What is anatomy? Anatomy includes those structures that can be seen grossly without the aid of magnification and microscopically with the aid of magnification. Typically, when used by itself, the term anatomy tends to mean gross or macroscopic anatomy, that is, the study of structures that can be seen without using a microscope. Microscopic anatomy, also called histology, is the study of cells and tissues using a microscope. Anatomy forms the basis for the practice of medicine. Anatomy leads the physician toward an understanding of a patient's disease, whether he or she is carrying out a physical examination or using the most advanced imaging techniques. Anatomy is also important for dentists, chiropractors, physical therapists, and all others involved in any aspect of patient treatment that begins with an analysis of clinical signs. The ability to interpret a clinical observation correctly is therefore the endpoint of a sound anatomical understanding. Observation and visualization are the primary techniques a student should use to learn anatomy. Anatomy is much more than just memorization of lists of names. Although the language of anatomy is important, the network of information needed to visualize the position of physical structures in a patient goes far beyond simple memorization. Knowing the names of the various branches of the external carotid artery is not the same as being able to visualize the course of the lingual artery from its origin in the neck to its termination in the tongue. Similarly, understanding the organization of the soft palate, how it is related to the oral and nasal cavities, and how it moves during swallowing is very different from being able to recite the names of its individual muscles and nerves. An understanding of anatomy requires an understanding of the context in which the terminology can be remembered. How can gross anatomy be studied? The term anatomy is derived from the Greek word temnein, meaning to cut. Clearly, therefore, the study of anatomy is linked at its root to dissection, although dissection of cadavers by students is now augmented, or even in some cases replaced, by viewing previously dissected material and plastic models, or using computer teaching modules and other learning aids. Anatomy can be studied following either a regional or a systemic approach. With a regional approach, each region of the body is studied separately, and all aspects of that region are studied at the same time. For example, if the thorax is to be studied, all of its structures are examined. This includes the vasculature, the nerves, the bones, the muscles, and all other structures and organs located in the region of the body defined as the thorax. After studying this region, the other regions of the body, i.e. the abdomen, pelvis, lower limb, upper limb, back, head, and neck, are studied in a similar fashion. In contrast, in a systemic approach, each system of the body is studied and followed throughout the entire body. For example, a study of the cardiovascular system looks at the heart and all of the blood vessels in the body. When this is completed, the nervous system, brain, spinal cord, and all the nerves might be examined in detail. This approach continues for the whole body until every system, including the nervous, skeletal, muscular, gastrointestinal, respiratory, lymphatic, and reproductive systems has been studied. Each of these approaches has benefits and deficiencies. The regional approach works very well if the anatomy course involves cadaver dissection, but falls short when it comes to understanding the continuity of an entire system throughout the body. Similarly, the systemic approach fosters an understanding of an entire system throughout the body, but it is very difficult to coordinate this directly with a cadaver dissection or to acquire sufficient detail. Important anatomical terms. The anatomical position. The anatomical position is the standard reference position of the body used to describe the location of structures. Figure 1.1. The body is in the anatomical position when standing upright with feet together, hands by the side, and face looking forward. The mouth is closed and the facial expression is neutral. The rim of bone under the eyes is in the same horizontal plane as the top of the opening to the ear, and the eyes are open and focused on something in the distance. The palms of the hands face forward with the fingers straight and together, and with the pad of the thumb turned 90 degrees to the pads of the fingers. The toes point forward, anatomical planes. Three major groups of planes pass through the body in the anatomical position. Figure 1.1. Figure 1.1. The anatomical position, planes in terms of location and orientation. The body. Coronal planes are oriented vertically and divide the body into anterior and posterior parts. And sagittal planes also are oriented vertically, but are at right angles to the coronal planes and divide the body into right and left parts. The plane that passes through the center of the body, dividing it into equal right and left halves, is termed the median sagittal plane. Transverse, horizontal, or axial planes divide the body into superior and inferior parts. Terms to describe location: anterior ventral and posterior dorsal, medial and lateral, superior and inferior. Three major pairs of terms are used to describe the location of structures relative to the body as a whole or to other structures. Figure 1.1. Anterior or ventral and posterior or dorsal describe the position of structures relative to the front and back of the body. For example, the nose is an anterior ventral structure, whereas the vertebral column is a posterior dorsal structure. Also, the nose is anterior to the ears, and the vertebral column is posterior to the sternum. Medial and lateral describe the position of structures relative to the median sagittal plane and the sides of the body. For example, the thumb is lateral to the little finger. The nose is in the median sagittal plane and is medial to the eyes, which are in turn medial to the external ears. Superior and inferior describe structures in reference to the vertical axis of the body. For example, the head is superior to the shoulders, and the knee joint is inferior to the hip joint. Proximal and distal, cranial and caudal, and rostral. Other terms used to describe positions include proximal and distal, cranial and caudal, and rostral. Proximal and distal are used with reference to being closer to or farther from a structure's origin, particularly in the limbs. For example, the hand is distal to the elbow joint. The glenohumeral joint is proximal to the elbow joint. These terms are also used to describe the relative positions of branches along the course of linear structures, such as airways, vessels, and nerves. For example, distal branches occur farther away toward the ends of the system, whereas proximal branches occur closer to and toward the origin of the system. Cranial toward the head and caudal toward the tail are sometimes used instead of superior and inferior, respectively. And rostral is used particularly in the head to describe the position of a structure with reference to the nose. For example, the forebrain is rostral to the hindbrain, superficial and deep. Two other terms used to describe the position of structures in the body are superficial and deep. These terms are used to describe the relative positions of two structures with respect to the surface of the body. For example, the sternum is superficial to the heart, and the stomach is deep to the abdominal wall. Superficial and deep can also be used in a more absolute fashion to define two major regions of the body. The superficial region of the body is external to the outer layer of deep fascia. Deep structures are enclosed by this layer. Structures in the superficial region of the body include the skin, superficial fascia, and mammary glands. Deep structures include most skeletal muscles and viscera. Superficial wounds are external to the outer layer of deep fascia, whereas deep wounds penetrate through it. Imaging, diagnostic imaging techniques. In 1895, Wilhelm Röntgen used the X-rays from a cathode ray tube to expose a photographic plate and produced the first radiographic exposure of his wife's hand. Over the past 35 years, there has been a revolution in body imaging, which has been paralleled by developments in computer technology, plain radiography. X-rays are photons, a type of electromagnetic radiation, and are generated from a complex X-ray tube, which is a type of cathode ray tube, figure 1.2. The X-rays are then collimated, i.e. directed through lead-lined shutters to stop them from fanning out to the appropriate area of the body. As the X-rays pass through the body, they are attenuated, reduced in energy by the tissues. Those X-rays that pass through the tissues interact with the photographic film in the body, and air attenuates X-rays a little, and fat attenuates X-rays more than air but water, and less than, when bone attenuates X-rays the most. These differences in attenuation result in differences in the level of exposure of the film. When the photographic film is developed, bone appears white on the film because this region of the film has been exposed to the least amount of X-rays. Air appears dark on the film because these regions were exposed to the greatest number of X-rays. Modifications to this X-ray technique allow a continuous stream of X-rays to be produced from the X-ray tube and collected on an input screen to allow real-time visualization of moving anatomical structures, barium studies, angiography, and fluoroscopy. Figure 1.3. Figure 1.2 cathode ray tube for the production of X-rays. Figure 1.3 fluoroscopy unit. Contrast agents. To demonstrate specific structures, such as bowel loops or arteries, it may be necessary to fill these structures with a substance that attenuates X-rays more than bowel loops or arteries do normally. It is, however, extremely important that these substances are non-toxic. Barium sulfate, an insoluble salt, is a non-toxic, relatively high-density agent that is extremely useful in the examination of the gastrointestinal tract. When a barium sulfate suspension is ingested, it attenuates X-rays and can therefore be used to demonstrate the bowel lumen. Figure 1.4. It is common to add air to the barium sulfate suspension by either ingesting fizzy granules or directly instilling air into the body cavity, as in a barium enema. This is known as a double contrast air-barium study. For some patients, it is necessary to inject contrast agents directly into arteries or veins. In this case, iodine-based molecules are suitable contrast agents. Iodine is chosen because it has a relatively high atomic mass and so markedly attenuates X-rays, but also, importantly, it is naturally excreted via the urinary system. Intraarterial and intravenous contrast agents are extremely safe and are well tolerated by most patients. Rarely, some patients have an anaphylactic reaction to intraarterial or intravenous injections, so the necessary precautions must be taken. Intraarterial and intravenous contrast agents not only help in visualizing the arteries and veins, but because they are excreted by the urinary system, can also be used to visualize the kidneys, ureter, and bladder in a process known as intravenous urography, subtraction angiography. During angiography, it is often difficult to appreciate the contrast agent in the vessels through the overlying bony structures. To circumvent this, the technique of subtraction angiography has been developed. Simply, one or two images are obtained before the injection of contrast media. These images are inverted such that a negative is created from the positive image. After injection of the contrast media into the vessels, a further series of images are obtained, demonstrating the passage of the contrast through the arteries into the veins and around the circulation. By adding the negative pre-contrast image to the positive post-contrast images, the bones and soft tissues are subtracted to produce a solitary image of contrast only. Before the advent of digital imaging, this was a challenge, but now the use of computers has made this technique relatively straightforward and instantaneous. Figure 1.5. 6-figure 1.4 barium sulfate follow-through. Figure 1.5 digital subtraction angiogram. Ultrasound. Ultrasonography of the body is widely used for all aspects of medicine. Ultrasound is a very high-frequency sound wave, not electromagnetic radiation, generated by piezoelectric materials such that a series of sound waves is produced. Importantly, the piezoelectric material can also receive the sound waves that bounce back from the internal organs. The sound waves are then interpreted by a powerful computer, and a real-time image is produced on the display panel. Developments in ultrasound technology, including the size of the probes and the frequency range, mean that a broad range of areas can now be scanned. Traditionally, ultrasound is used for assessing the abdomen, figure 1.6, and the fetus in pregnant women. Ultrasound is also widely used to assess the eyes, neck, soft tissues, and peripheral musculoskeletal system. Probes have been placed on endoscopes, and endoluminal ultrasound of the esophagus, stomach, and duodenum is now routine. Endocavity ultrasound is carried out most commonly to assess the genital tract in women using a transvaginal or transrectal route. In men, transrectal ultrasound is the imaging method of choice to assess the prostate in those with suspected prostate hypertrophy or malignancy. Doppler ultrasound. Doppler ultrasound enables determination of flow, its direction, and its velocity within a vessel using simple ultrasound techniques. Sound waves bounce off moving structures and are returned. The degree of frequency shift determines whether the object is moving away from or toward the probe and the speed at which it is traveling. Precise measurements of blood flow and blood velocity can therefore be obtained, which in turn can indicate sites of blockage in blood vessels. Computed tomography. Computed tomography CT was invented in the 1970s by Sir Godfrey Hounsfield, who was awarded the Nobel Prize in Medicine in 1979. Since this inspired invention, there have been many generations of CT scanners. A CT scanner obtains a series of images of the body slices in the axial plane. The patient lies on a bed, an X-ray tube passes around the body, figure 1.7, and a series of images are obtained. A computer carries out a complex mathematical transformation on the multitude of images to produce the final image, figure 1.8. Magnetic resonance imaging. Nuclear magnetic resonance imaging was first described in 1946 and used to determine the structure of complex. Figure 1.6 ultrasound examination of the abdomen. Figure 1.7 computed tomography scanner. Molecules. The process of magnetic resonance imaging MRI is dependent on the free protons in the hydrogen nuclei in molecules of water, H2O. Because water is present in almost all biological tissues, the hydrogen proton is ideal. The protons within a patient's hydrogen nuclei can be regarded as small bar magnets which are randomly oriented in space. The patient is placed in a strong magnetic field which aligns the bar magnets. When a pulse of radio waves is passed through the patient, the magnets are deflected, and as they return to their aligned position, they emit small radio pulses. The strength and frequency of the emitted pulses and the time it takes for the protons to return to their pre-excited state produce a signal. These signals are analyzed by a powerful computer and an image is created, figure 1.9. By altering the sequence of pulses to which the protons are subjected, different properties of the protons can be assessed. These properties are referred to as the weighting of the scan. By altering the pulse sequence and the scanning parameters, T1 weighted images figure 1.10a and T2 weighted images figure 1.10b can be obtained. These two types of imaging sequences provide differences in image contrast, which accentuate and optimize different tissue characteristics. From the clinical point of view, one-weighted images show dark fluid and bright fat. For example, within the brain, the cerebrospinal fluid, CSF, is dark. T2-weighted images demonstrate a bright signal from fluid and an intermediate signal from fat. For example, in the brain, the CSF appears white. MRI can also be used to assess flow within vessels and to produce complex angiograms of the peripheral and cerebral circulation. Diffusion-weighted imaging. Diffusion-weighted imaging provides information on the degree of Brownian motion of water molecules in various tissues. There is relatively free diffusion in extracellular spaces and more restricted diffusion in intracellular spaces. In tumors and infarcted tissue, there is an increase in intracellular fluid water molecules compared with the extracellular fluid environment, resulting in overall increased restricted diffusion, and therefore identification of abnormal from normal tissue. Nuclear medicine imaging. Nuclear medicine involves imaging using gamma rays, which are another type of electromagnetic radiation. Figure 1.8, computed tomography scan of the abdomen at vertebral level L2. Figure 1.9, attenuated Mr. image in the sagittal plane of the pelvic viscera in a woman. The important difference between gamma rays and X-rays is that gamma rays are produced from within the nucleus of an atom when an unstable nucleus decays, whereas X-rays are produced by bombarding an atom with electrons. For an area to be visualized, the patient must receive a gamma ray emitter, which must have a number of properties to be useful, including a reasonable half-life, e.g. 6 to 24 hours, an easily measurable gamma ray, and figure 1.1t, 1-weighted A and T2 weighted B, Mr. images of the brain in the coronal plane, energy deposition in as low a dose as possible in the patient's tissues. The most commonly used radionuclide radioisotope is technetium-99m. This may be injected as a technetium salt or combined with other complex molecules, for example by combining technetium-99m with methylene diphosphonate MDP, a radiopharmaceutical is produced. When injected into the body, this radiopharmaceutical specifically binds to bone, allowing assessment of the skeleton. Similarly, combining technetium-9m with other compounds permits assessment of other parts of the body, for example, the urinary tract and cerebral blood flow. Depending on how the radiopharmaceutical is absorbed, distributed, metabolized, and excreted by the body after injection, images are obtained using a gamma camera, figure 1.11, positron emission tomography. Positron emission tomography, PET, is an imaging modality for detecting positron-emitting radionuclides. A positron is an anti-electron, which is a positively charged particle of antimatter. Positrons are emitted from the decay of proton-rich radionuclides. Most of these radionuclides are made in a cyclotron and have extremely short half-lives. The most commonly used PET radionuclide is fluorodeoxyglucose FDG, labeled with fluorine 18, a positron. Figure 1.11, a gamma camera emitter. Tissues that are actively metabolizing glucose take up this compound, and the resulting localized high concentration of this molecule compared to background emission is detected as a hot spot. PET has become an important imaging modality in the detection of cancer and the assessment of its treatment and recurrence. Single photon emission computed tomography. Single photon emission computed tomography SPECT is an imaging modality for detecting gamma rays emitted from the decay of injected radionuclides such as technetium-99m, iodine-123, or iodine-131. The rays are detected by a 360-degree rotating camera, which allows the construction of 3D images. SPECT can be used to diagnose a wide range of disease conditions, such as coronary artery disease and bone fractures. Image interpretation. Imaging is necessary in most clinical specialties to diagnose pathological changes to tissues. It is paramount to appreciate what is normal and what is abnormal, an appreciation of how the image is obtained, what the normal variations are, and what technical considerations are necessary to obtain a radiological diagnosis. Without understanding the anatomy of the region imaged, it is impossible to comment on the abnormal. Plain radiography. Plain radiographs are undoubtedly the most common form of image obtained in a hospital or local practice. Before interpretation, it is important to know about the imaging technique and the views obtained as standard. In most instances, apart from chest radiography, the X-ray tube is 1 minute away from the X-ray film. The object in question, for example, a hand or a foot, is placed upon the film. When describing subject placement for radiography, the part closest to the X-ray tube is referred to first, and that closest to the film is referred to second. For example, when positioning a patient for an anterior-posterior AP radiograph, the more anterior part of the body is closest to the tube, and the posterior part is closest to the film. When X-rays are viewed on a viewing box, the right side of the patient is placed to the observer's left. Therefore, the observer views the radiograph as though looking at a patient in the anatomical position, or chest radiograph. The chest radiograph is one of the most commonly requested plain radiographs. An image is taken with the patient erect and placed posterior-anteriorly PA chest. Radiograph, that is, with the patient's back closest to the X-ray tube. Occasionally, when patients are too unwell to stand erect, films are obtained on the bed in an anteroposterior AP position. These films are less standardized than PA films, and caution should always be taken when interpreting AP radiographs. The plain chest radiograph should always be checked for quality. Film markers should be placed on the appropriate side. Occasionally, patients have dextrocardia, which may be misinterpreted if the film marker is placed inappropriately. A good quality chest radiograph will demonstrate the lungs, cardiomediastinal contour, diaphragm, ribs, and peripheral soft tissues. Abdominal radiograph. Plain abdominal radiographs are obtained in the AP supine position. From time to time, an erect plain abdominal radiograph is obtained when small bowel obstruction is suspected. Gastrointestinal contrast examinations. High-density contrast medium is ingested to opacify the esophagus, stomach, small bowel, and large bowel. As described previously, P6, the bowel is insufflated with air or carbon dioxide to provide a double contrast study. In many countries, endoscopy has superseded upper gastrointestinal imaging, but the mainstay of imaging the large bowel is the double contrast barium enema. Typically, the patient needs to undergo bowel preparation, in which powerful cathartics are used to empty the bowel. At the time of the examination, a small tube is placed into the rectum and a barium suspension is run into the large bowel. The patient undergoes a series of twists and turns so that the contrast passes through the entire large bowel. The contrast is emptied, and air is passed through the same tube to insufflate the large bowel. A thin layer of barium coats the normal mucosa, allowing mucosal detail to be visualized. See Figure 1.4. Urological contrast studies. Intravenous urography is the standard investigation for assessing the urinary tract. Intravenous contrast medium is injected, and images are obtained as the medium is excreted through the kidneys. A series of films are obtained during this period, from immediately after the injection up to approximately 20 minutes later, when the bladder is full of contrast medium. This series of radiographs demonstrates the kidneys, ureters, and bladder, and enables assessment of the retroperitoneum and other structures that may press on the urinary tract. Computed tomography. Computed tomography is the preferred terminology rather than computerized tomography, though both terms are used interchangeably by physicians. It is important for the student to understand the presentation of images. Most images are acquired in the axial plane and viewed such that the observer looks from below and upward toward the head from the foot of the bed. By implication, the right side of the patient is on the left side of the image end. The uppermost border of the image is anterior. Many patients are given oral and intravenous contrast media to differentiate bowel loops from other abdominal organs and to assess the vascularity of normal anatomical structures. When intravenous contrast is given, the earlier the images are obtained, the greater the likelihood of arterial enhancement. As the time is delayed between injection and image acquisition, a venous phase and an equilibrium phase are also obtained. The great advantage of CT scanning is the ability to extend and compress the grayscale to visualize the bones, soft tissues, and visceral organs. Altering the window settings and window centering provides the physician with specific information about these structures. Magnetic resonance imaging. There is no doubt that MRI has revolutionized the understanding and interpretation of the brain and its coverings. Furthermore, it has significantly altered the practice of musculoskeletal medicine and surgery. Images can be obtained in any plane and in most sequences. Typically, the images are viewed using the same principles as CT. Intravenous contrast agents are also used to further enhance tissue contrast. Typically, MRI contrast agents contain paramagnetic substances, e.g., gadolinium and manganese. Nuclear medicine imaging. Most nuclear medicine images are functional studies. Images are usually interpreted directly from a computer, and a series of representative films are obtained for clinical use, safety, and imaging. Whenever a patient undergoes an X-ray or nuclear medicine investigation, a dose of radiation is given, Table 1.1. As a general principle, it is expected that the dose given is as low as reasonably possible for a diagnostic image to be obtained. Numerous laws govern the amount of radiation exposure that a patient can undergo for a variety of procedures, and these are monitored to prevent any excess or additional dosage. Whenever a radiograph is booked, the clinician ordering the procedure must appreciate its necessity and understand the dose given to the patient to ensure that the benefits significantly outweigh the risks. Imaging modalities such as ultrasound and MRI are ideal because they do not impart significant risk to the patient. Moreover, ultrasound imaging is the modality of choice for assessing the fetus. Any imaging device is expensive, and consequently, the more complex the imaging technique, e.g. MRI, the more expensive the investigation. Investigations must be carried out judiciously, based on a sound clinical history and examination, for which an understanding of anatomy is vital. Table 1.1. The approximate dosage of radiation exposure as an order of magnitude, typical equivalent duration effective of background examination dose, MSV exposure chest radiograph 0.02. 3 days abdomen 1, 6 months intravenous urography 2.50, 14 months CT scan of head 2.30, 1 year. CT scan of abdomen 10, 4 5 years, and pelvis. Body systems. Skeletal system. The skeleton can be divided into two subgroups: the axial skeleton and the appendicular skeleton. The axial skeleton consists of the bones of the skull, cranium, vertebral column, ribs, and sternum, whereas the appendicular skeleton consists of the bones of the upper and lower limbs, figure 1.12. The skeletal system consists of cartilage and bone. Cartilage. Cartilage is an avascular form of connective tissue consisting of extracellular fibers embedded in a matrix that contains cells localized in small cavities. The amount and kind of extracellular fibers in the matrix varies depending on the type of cartilage. In heavy weight-bearing areas or areas prone to pulling forces, the amount of collagen is greatly increased and the cartilage is almost inextensible. In contrast, in areas where weight-bearing demands and stress are less, cartilage containing elastic fibers and fewer collagen fibers is common. The functions of cartilage are to support soft tissues, provide a smooth gliding surface for bone articulations at joints, and enable the development and growth of long bones. There are 3 types of cartilage. Hyaline. Most common matrix contains a moderate amount of collagen fibers, e.g. articular surfaces of bones is elastic. Matrix contains collagen fibers along with a large number of elastic fibers, e.g. external ear. And fibrocartilage. Matrix contains a limited number of cells and ground substance amidst a substantial amount of collagen fibers, e.g. intervertebral discs. Cartilage is nourished by diffusion and has no blood vessels, lymphatics, or nerves. Bone. Bone is a calcified, living connective tissue that forms the majority of the skeleton. It consists of an intercellular calcified matrix, which also contains collagen fibers, and several types of cells within the matrix. Bones function as supportive structures for the body, protectors of vital organs. It sends reservoirs of calcium and phosphorus, and levers on which muscles act to produce movement, and containers for blood-producing cells. There are 2 types of bone, compact and spongy, trabecular or cancellous. Compact bone is dense bone that forms the outer shell of all bones and surrounds spongy bone. Spongy bone consists of spicules of bone enclosing cavities containing blood-forming cells, marrow. Classification of bones is by shape. Long bones are tubular, e.g. humerus and upper limb, femur and lower limb. And short bones are cuboidal, e.g. bones of the wrist and ankle. Wing and flat bones consist of 2 compact bone plates separated by spongy bone, e.g. skull. Irregular bones are bones with various shapes, e.g. bones of the face. Sesamoid bones are round or oval bones that develop in tendons. In the clinic, accessory and sesamoid bones. These are extra bones that are not usually found as part of the normal skeleton, but can exist as a normal variant in many people. They are typically found in multiple locations in the wrist and hands, ankles, and feet. Figure 1.13. These should not be mistaken for fractures. On imaging, sesamoid bones are embedded within tendons, the largest of which is the patella. There are many other sesamoids in the body, particularly in tendons of the hands and feet, and most frequently in flexor tendons of the thumb and big toe. Degenerative and inflammatory changes of, as well as mechanical stresses on, the accessory bones and sesamoids can cause pain, which can be treated with physiotherapy and targeted steroid injections, but in some severe cases it may be necessary to surgically remove the bone. Figure 1.1, 3 accessory and sesamoid bones. A radiograph of the ankle region showing an accessory bone, ostrigonum. B radiograph of the feet showing numerous sesamoid bones and an accessory bone, os navicular. Bones are vascular and are innervated. Generally, an adjacent artery gives off a nutrient artery, usually one per bone, that directly enters the internal cavity of the bone and supplies the marrow, spongy bone, and inner layers of compact bone. In addition, all bones are covered externally, except in the area of a joint where articular cartilage is present, by a fibrous connective tissue membrane called the periosteum, which has the unique capability of forming new bone. This membrane receives blood vessels whose branches supply the outer layers of compact bone. A bone stripped of its periosteum will not survive. Nerves accompany the clinic determination of skeletal age. Throughout life, the bones develop in a predictable way to form the skeletally mature adult at the end of puberty. In Western countries, skeletal maturity tends to occur between the ages of 20 and 25 years. However, this may well vary according to geography and socioeconomic conditions. Skeletal maturity will also be determined by genetic factors and disease states. Up until the age of skeletal maturity, bony growth and development follows a typically predictable ordered state, which can be measured through either ultrasound, plain radiographs, or MRI scanning. Typically, the non-dominant left hand is radiographed, and the radiograph is compared to a series of standard radiographs. From these images, the bone age can be determined, figure 1.14, in certain disease states, such as malnutrition and hypothyroidism. Bony maturity may be slow. If the skeletal bone age is significantly reduced from the patient's true age, treatment may be required. In the healthy individual, the bone age accurately represents the true age of the patient. This is important in determining the true age of the subject. This may also have medico-legal importance. Vessels that supply the bone and the periosteum. Most of the nerves passing into the internal cavity with the nutrient artery are vasomotor fibers that regulate blood flow. Bone itself has few sensory nerve fibers. On the other hand, the periosteum is supplied with numerous sensory nerve fibers and is very sensitive to any type of injury. Developmentally, all bones come from mesenchyme by either intramembranous ossification, in which mesenchymal models of bones undergo ossification, or endochondral ossification, in which cartilaginous models of bones form from mesenchyme and undergo ossification. Figure 1.14. A developmental series of radiographs showing the progressive ossification of carpal wrist bones from 3A to 10D years of age. Clinic, bone marrow transplants. But bone marrow serves an important function. There are two types of bone marrow: red marrow, otherwise known as myeloid tissue, and yellow marrow. Red blood cells, platelets, and most white blood cells arise from within the red marrow. In the yellow marrow, a few white cells are made. However, this marrow is dominated by large fat globules, producing its yellow appearance. Figure 1.15. From birth, most of the body's marrow is red. However, as the subject ages, more red marrow is converted into yellow marrow within the medulla of the long and flat bones. Bone marrow contains two types of stem cells. Hemopoietic stem cells give rise to the white blood cells, red blood cells, and platelets. Mesenchymal stem cells differentiate into structures that form bone, cartilage, and muscle. There are a number of diseases that may involve the bone marrow, including infection and malignancy, in patients who develop a bone marrow malignancy, e.g. leukemia. It may be possible to harvest non-malignant cells from the patient's bone marrow or cells from another person's bone marrow. The patient's own marrow can be destroyed with chemotherapy or radiation, and the new cells infused. This treatment is bone marrow transplantation, figure 1.15t. One weighted image in the coronal plane demonstrating the relatively high signal intensity returned from the femoral heads and proximal femoral necks, consistent with yellow marrow. In this young patient, the vertebral bodies return an intermediate darker signal that represents red marrow. There is relatively little fat in these vertebrae, hence the lower signal return. Clinic: bone fractures. Fractures occur in normal bone because of abnormal load or stress in which the bone gives way, figure 1.16a. Fractures may also occur in bone that is of poor quality osteoporosis. In such cases, a normal stress is placed upon a bone that is not of sufficient quality to withstand this force and subsequently fractures. In children whose bones are still developing, fractures may occur across the growth plate or across the shaft. These shaft fractures typically involve partial cortical disruption, similar to breaking a branch of a young tree, hence they are termed green stick fractures. After a fracture has occurred, the natural response is to heal the fracture. Between the fracture margins, a blood clot is formed into which new vessels grow. A jelly-like matrix is formed, and further migration of collagen-producing cells occurs. On this soft tissue framework, calcium hydroxyapatite is produced by osteoblasts and forms insoluble crystals, and then bone matrix is laid down. As more bone is produced, a callus can be demonstrated forming across the fracture site. Treatment of fractures requires a fracture line reduction. If this cannot be maintained in a plaster of Paris cast, it may require internal or external fixation with screws and metal rods, figure 1.16b. A vascular necrosis. In the clinic, figure 1.16 radiograph lateral view showing fracture of the ulna at the elbow joint A and repair of this fracture B using internal fixation with a plate and multiple screws. A vascular necrosis is cellular death of bone resulting from a temporary or permanent loss of blood supply to that bone. A vascular necrosis may occur in a variety of medical conditions, some of which have an etiology that is less than clear. A typical site for a vascular necrosis is a fracture across the femoral neck in an elderly patient. In these patients, there is loss of continuity of the cortical medullary blood flow, with loss of blood flow deep to the retinacular fibers. This essentially renders the femoral head bloodless. It subsequently undergoes necrosis and collapses, figure 1.17. In these patients, it is necessary to replace the femoral head with a prosthesis, figure 1.17 image of the hip joints demonstrating loss of height of the right femoral head with juxta-articular bony sclerosis and subchondral cyst formation secondary to a vascular necrosis. There is also significant wasting of the muscle supporting the hip, which is secondary to disuse and pain. In the clinic, epiphyseal fractures. As the skeleton develops, there are stages of intense growth typically around the ages of 7 to 10 years and later in puberty. These growth spurts are associated with increased cellular activity around the growth plate between the head and shaft of a bone. This increase in activity renders the growth plates more vulnerable to injuries, which may occur from dislocation across a growth plate or fracture through a growth plate. Occasionally, an injury may result in growth plate compression, destroying that region of the growth plate, which may result in asymmetrical growth across that joint region. All fractures across the growth plate must be treated with care and expediency, requiring fracture reduction. Joints. The sites where two skeletal elements come together are termed joints. The two general categories of joints, figure 1.18, are those in which the skeletal elements are separated by a cavity, i.e., synovial joints, and there is no cavity and the components are held together by connective tissue, i.e., solid joints. Blood vessels that cross over a joint and nerves that innervate muscles acting on a joint usually contribute articular branches to that joint. Synovial joints. Synovial joints are connections between skeletal components where the elements involved are separated by a narrow articular cavity, figure 1.19. In addition to containing an articular cavity, these joints have a number of characteristic features. First, a layer of cartilage, usually hyaline cartilage, covers the articulating surfaces of the skeletal elements. In other words, bony surfaces do not normally contact one another directly. As a consequence, when these joints are viewed in normal radiographs, a wide gap seems to separate the adjacent bones because the cartilage that covers the articulating surfaces is more transparent to X-rays than bone. A second characteristic feature of synovial joints is the presence of a joint capsule consisting of an inner synovial membrane and an outer fibrous membrane. Figure 1.18 joints, A. Synovial joint, B. Solid joint. So the synovial membrane attaches to the margins of the joint surfaces at the interface between the cartilage and bone and encloses the articular cavity. The synovial membrane is highly vascular and produces synovial fluid, which percolates into the articular cavity and lubricates the articulating surfaces. Closed sacs of synovial membrane also occur outside joints, where they form synovial bursae or tendon sheaths. Bursae often intervene between structures, such as tendons and bone, tendons and joints, or skin and bone, and reduce the friction of one structure moving over the other. Tendon sheaths surround tendons and also reduce friction. The fibrous membrane is formed by dense connective tissue and surrounds and stabilizes the joint. Parts of the fibrous membrane may thicken to form ligaments, which further stabilize the joint. Ligaments outside the capsule usually provide additional reinforcement. Another common but not universal feature of synovial joints is the presence of additional structures within the area enclosed by the capsule or synovial membrane, such as articular discs, usually composed of fibrocartilage, fat pads, and tendons. Articular discs absorb compression forces, adjust to changes in the contours of joint surfaces during movements, and increase the range of movements that can occur at joints. Fat pads usually occur between the synovial membrane and the capsule and move into and out of regions as joint contours change during movement. Redundant regions of the synovial membrane and fibrous membrane allow for large movements at joints. Descriptions of synovial joints based on shape and movement. Synovial joints are described based on shape and movement. Based on the shape of their articular surfaces, synovial joints are described as plane, flat, hinge, pivot, bicondylar, two sets of contact points, condylar, ellipsoid, saddle, and ball and socket. Based on movement, synovial joints are described as uniaxial movement in one plane, biaxial movement in two planes, and multiaxial movement in three planes. Hinge joints are uniaxial, whereas ball and socket joints are multiaxial. Specific types of synovial joints. Figure 1.20, plane joints, allow sliding or gliding movements when one bone moves across the surface of another, e.g. acromioclavicular joint. Hinge joints allow movement around one axis that passes transversely through the joint, permit flexion and extension, e.g. elbow humeral ulnar joint. Pivot joints allow movement around one axis that passes longitudinally along the shaft of the bone, permit rotation, e.g. atlantoaxial joint. Bicondylar joints allow movement mostly in one axis with limited rotation around a second axis, formed by two convex condyles that articulate with concave or flat surfaces, e.g. knee joint. Condylar ellipsoid joints allow movement around two axes that are at right angles to each other, permit flexion, extension, abduction, adduction, and circumduction limited, e.g. wrist joint. And saddle joints allow movement around two axes that are at right angles to each other. The articular surfaces are saddle, shaped, permit flexion, extension, abduction, adduction, and circumduction, e.g., carpometacarpal joint of the thumb, wall and socket joints. Allow movement around multiple axes, permit flexion, extension, abduction, adduction, circumduction, and rotation, e.g., hip joint, solid joints. Solid joints are connections between skeletal elements where the adjacent surfaces are linked together either by fibrous connective tissue or by cartilage, usually fibrocartilage. Figure 1.21. Movements at these joints are more restricted than at synovial joints. Fibrous joints include sutures, gomphoses, and syndesmoses, and sutures occur only in the skull where adjacent bones are linked by a thin layer of connective tissue termed a sutural ligament. Gomphoses occur only between the teeth and adjacent bone. In these joints, short collagen tissue fibers in the periodontal ligament run between the root of the tooth and the bony socket. And syndesmoses are joints in which two adjacent bones are linked by a ligament. Examples are the ligamentum flavum, which connects adjacent vertebra laminae, and an interosseous membrane, which links, for example, the radius and ulna in the forearm. Cartilaginous joints include synchondroses and symphyses. Figure 1.20 various types of synovial joints. A. Condylar wrist. B. Gliding radioulnar. C. Hinge elbow. D. Ball and socket hip. E. Saddle carpometacarpal of thumb. F. Pivot atlantoaxial. Figure 1.21 solid joints. Synchondroses occur where two ossification centers in a developing bone remain separated by a layer of cartilage. For example, the growth plate that occurs between the head and shaft of developing long bones. These joints allow bone growth and eventually become completely ossified. And symphyses occur where two separate bones are interconnected by cartilage. Most of these types of joints occur in the midline and include the pubic symphysis between the two pelvic bones and intervertebral discs between adjacent vertebrae. Clinic: degenerative joint disease. Degenerative joint disease is commonly known as osteoarthritis or osteoarthrosis. The disorder is related to aging but not caused by aging. Typically, there are decreases in water and proteoglycan content within the cartilage. The cartilage becomes more fragile and more susceptible to mechanical disruption. Figure 1.22. As the cartilage wears, the underlying bone becomes fissured and also thickens. Synovial fluid may be forced into small cracks that appear in the bone's surface, which produces large cysts. Furthermore, reactive juxtaarticular bony nodules are formed, osteophytes, figure 1.23. As these processes occur, there is slight deformation which alters the biomechanical forces through the joint. This in turn creates abnormal stresses, which further disrupt the joint. Figure 1.22. This operative photograph demonstrates the focal areas of cartilage loss in the patella and femoral condyles throughout the knee joint. In the United States, osteoarthritis accounts for up to 1/4 of primary healthcare visits and is regarded as a significant problem. The etiology of osteoarthritis is not clear. However, osteoarthritis can occur secondary to other joint diseases, such as rheumatoid arthritis and infection. Overuse of joints and abnormal strains, such as those experienced by people who play sports, often cause one to be more susceptible to chronic joint osteoarthritis. Various treatments are available, including weight reduction, proper exercise, anti-inflammatory drug treatment, and joint replacement. Figure 1.24. Figure 1.23. This radiograph demonstrates the loss of joint space in the medial compartment and presence of small spiky osteophytic regions at the medial lateral aspect of the joint. In the clinic, Cond, figure 1.24 after knee replacement. This radiograph shows the position of the prosthesis. In the clinic, joint replacement. Joint replacement is undertaken for a variety of reasons. These predominantly include degenerative joint disease and joint destruction. Joints that have severely degenerated or lack their normal function are painful. In some patients, the pain may be so severe that it prevents them from leaving the house and undertaking even the smallest of activities without discomfort. Large joints are commonly affected, including the hip, knee, and shoulder. However, with ongoing developments in joint replacement materials and surgical techniques, even small joints of the fingers can be replaced. Typically, both sides of the joint are replaced. In the hip joint, the acetabulum will be reamed, and a plastic or metal cup will be introduced. The femoral component will be fitted precisely to the femur and cemented in place. Figure 1.25. Most patients derive significant benefit from joint replacement and continue to lead an active life afterward. In a minority of patients who have been fitted with a metal acetabular cup and metal femoral component, an aseptic lymphocyte-dominated vasculitis associated lesion alveol may develop, possibly caused by a hypersensitivity response to the release of metal ions in adjacent tissues. These patients often have chronic pain and might need additional surgery to replace these joint replacements with safer models. Arthroscopy. Arthroscopy is a technique of visualizing the inside of a joint using a small telescope placed through a tiny incision in the skin. Arthroscopy can be performed in most joints. However, it is most commonly performed in the knee, shoulder, ankle, and hip joints. Arthroscopy allows the surgeon to view the inside of the joint and its contents. Notably, in the knee, the menisci and the ligaments are easily seen, and it is possible using separate puncture sites and specific instruments to remove the menisci and replace the cruciate ligaments. The advantages of arthroscopy are that it is performed through small incisions. It enables patients to quickly recover and return to normal activity, and it only requires either a light anesthetic or regional anesthesia during the procedure. Figure 1.25. This is a radiograph, anterior-posterior view of the pelvis after a right total hip replacement. There are additional significant degenerative changes in the left hip joint, which will also need to be replaced. Skin and fascias. Skin. The skin is the largest organ of the body. It consists of the epidermis and the dermis. The epidermis is the outer cellular layer of stratified squamous epithelium, which is vascular and varies in thickness. The dermis is a dense bed of vascular connective tissue. The skin functions as a mechanical and permeability barrier and as a sensory and thermoregulatory organ. It also can initiate primary immune responses. Fascia. Fascia is connective tissue containing varying amounts of fat that separate, support, and interconnect organs and structures, enable movement of one structure relative to another, and allow the transit of vessels and nerves from one area to another. There are two general categories of fascia, superficial and deep, and superficial subcutaneous fascia lies just deep to and is attached to the dermis of the skin. It is made up of loose connective tissue, usually containing a large amount of fat. The thickness of the superficial fascia subcutaneous tissue varies considerably, both from one area of the body to another and from one individual to another. The superficial fascia allows movement of the skin over deeper areas of the body, acts as a conduit for vessels and nerves coursing to and from the skin, and serves as an energy fat reservoir. Deep fascia usually consists of dense, organized connective tissue. The outer layer of deep fascia is attached to the deep surface of the superficial fascia and forms a thin fibrous covering over most of the deeper region of the body. Inward extensions of this fascial layer form intermuscular septa that compartmentalize groups of muscles with similar functions and innervations. Other extensions surround individual muscles and groups of vessels and nerves, forming an investing fascia. Near some joints, the deep fascia thickens, forming retinacula. These fascial retinacula hold tendons in place and prevent them from bowing during movements at the joints. Finally, there is a layer of deep fascia separating the membrane lining the abdominal cavity, the parietal peritoneum, from the fascia covering the deep surface of the muscles of the abdominal wall, the transversalis fascia. This layer is referred to as extraperitoneal fascia. A similar layer of fascia in the thorax is termed the endothoracic fascia. In the clinic, the importance of fascias. A fascia is a thin band of tissue that surrounds muscles, bones, organs, nerves, and blood vessels, and often remains uninterrupted as a 3D structure between tissues. It provides important support for tissues and can provide a boundary between structures. Clinically, fascias are extremely important because they often limit the spread of infection and malignant disease. When infections or malignant diseases cross a fascial plane, a primary surgical clearance may require a far more extensive dissection to render the area free of tumor or infection. A typical example of the clinical importance of a fascial layer would be of that covering the psoas muscle. Infection within an intervertebral body secondary to tuberculosis can pass laterally into the psoas muscle. Pus fills the psoas muscle but is limited from further spread by the psoas fascia, which surrounds the muscle and extends inferiorly into the groin, pointing below the inguinal ligament. Clinic: placement of skin incisions and scarring. Surgical skin incisions are ideally placed along or parallel to Langer's lines, which are lines of skin tension that correspond to the orientation of the dermal collagen fibers. They tend to run in the same direction as the underlying muscle fibers, and incisions that are made along these lines tend to heal better with less scarring. In contrast, incisions made perpendicular to Langer's lines are more likely to heal with a prominent scar, and in some severe cases can lead to raised, firm, hypertrophic, or keloid scars. Muscular system. The muscular system is generally regarded as consisting of one type of muscle found in the body, skeletal muscle. However, there are two other types of muscle tissue found in the body, smooth muscle and cardiac muscle, that are important components of other systems. These three types of muscle can be characterized by whether they are controlled voluntarily or involuntarily, whether they appear striated, striped, or smooth, and whether they are associated with the body wall somatic or with organs and blood vessels visceral. Skeletal muscle forms the majority of the muscle tissue in the body. It consists of parallel bundles of long, multinucleated fibers with transverse stripes, is capable of powerful contractions, and is innervated by somatic and branchial motor nerves. This muscle is used to move bones and other structures and provides support and gives form to the body. Individual skeletal muscles are often named on the basis of shape, e.g. rhomboid major muscle, attachments, e.g. sternohyoid muscle function, e.g. flexor pollicis, longest muscle, position, e.g. palmar interosseous muscle, or fiber orientation, e.g. external oblique muscle, and cardiac muscle is striated muscle found only in the walls of the heart, myocardium, and in some of the large vessels close to where they join the heart. It consists of a branching network of individual cells linked electrically and mechanically to work as a unit. Its contractions are less powerful than those of skeletal muscle, and it is resistant to fatigue. Cardiac muscle is innervated by visceral motor nerves. In smooth muscle, absence of stripes consists of elongated or spindle-shaped fibers capable of slow and sustained contractions. It is found in the walls of blood vessels tunica media, associated with hair follicles in the skin, located in the eyeball, and found in the walls of various structures associated with the gastrointestinal, respiratory, genitourinary, and urogenital systems. Smooth muscle is innervated by visceral motor nerves. In the clinic, muscle injuries and strains. Muscle injuries and strains tend to occur in specific muscle groups and usually are related to a sudden exertion and muscle disruption. They typically occur in athletes. Muscle tears may involve a small interstitial injury up to a complete muscle disruption. Figure 1.26. It is important to Figure 1.2. Axial inversion recovery MCAR imaging series, which suppresses fat and soft tissue and leaves high signal intensity where fluid is seen. A muscle tear in the right adductor longus with edema in and around the muscle is shown. In the clinic, muscle paralysis. Muscle paralysis is the inability to move a specific muscle or muscle group and may be associated with other neurological abnormalities, including loss of sensation. Major causes include stroke, trauma, poliomyelitis, and iatrogenic factors. Paralysis may be due to abnormalities in the brain, the spinal cord, and the nerves supplying the muscles. In the long term, muscle paralysis will produce secondary muscle wasting and overall atrophy of the region due to disuse. In the clinic, muscle atrophy is a wasting disorder of muscle. It can be produced by a variety of causes, which include nerve damage to the muscle and disuse. Muscle atrophy is an important problem in patients who have undergone long-term rest or disuse, requiring extensive rehabilitation and muscle-building exercises to maintain normal activities of daily living, identify which muscle groups are affected, and the extent of the tear to facilitate treatment and obtain a prognosis, which will determine the length of rehabilitation necessary to return to normal activity. Cardiovascular system. The cardiovascular system consists of the heart, which pumps blood throughout the body, and the blood vessels, which are a closed network of tubes that transport the blood. There are 3 types of blood vessels: arteries, which transport blood away from the heart, and veins, which transport blood toward the heart. Capillaries, which connect the arteries and veins, are the smallest of the blood vessels and are where oxygen, nutrients, and waste are exchanged within the tissues. The walls of the blood vessels of the cardiovascular system usually consist of 3 layers or tunics: tunica externa adventitia, the outer connective tissue layer; tunica media, the middle smooth muscle layer, may also contain varying amounts of elastic fibers in medium and large arteries; and tunica intima, the inner endothelial lining of the blood vessels. Arteries are usually further subdivided into 3 classes, according to the variable amounts of smooth muscle and elastic fibers contributing to the thickness of the tunica media, the overall size of the vessel, and its function. Large elastic arteries contain substantial amounts of elastic fibers in the tunica media, allowing expansion and recoil during the normal cardiac cycle. This helps maintain a constant flow of blood during diastole. Examples of large elastic arteries are the aorta, the brachiocephalic trunk, the left common carotid artery, the left subclavian artery, and the pulmonary trunk. Medium muscular arteries are composed of a tunica media that contains mostly smooth muscle fibers. This characteristic allows these vessels to regulate their diameter and control the flow of blood to different parts of the body. Examples of medium muscular arteries are most of the named arteries, including the femoral, axillary, and radial arteries. And small arteries and arterioles control the filling of the capillaries and directly contribute to the arterial pressure in the vascular system. Veins also are subdivided into 3 classes. Large veins contain some smooth muscle in the tunica media, but the thickest layer is the tunica externa. Examples of large veins are the superior vena cava, the inferior vena cava, and the portal vein. And small and medium veins contain small amounts of smooth muscle, and the thickest layer is the tunica externa. Examples of small and medium veins are superficial veins in the upper and lower limbs and deeper veins of the leg and forearm. Unvenules are the smallest veins and drain the capillaries. Although veins are similar in general structure to arteries, they have a number of distinguishing features, and the walls of veins, specifically the tunica media, are thin. The luminal diameters of veins are large. There often are multiple veins, venae comitantes, closely associated with arteries in peripheral regions. And valves often are present in veins, particularly in peripheral vessels inferior to the level of the heart. These are usually paired cusps that facilitate blood flow toward the heart. More specific information about the cardiovascular system and how it relates to the circulation of blood throughout the body will be discussed where appropriate in each of the succeeding chapters of the text. Clinic. Atherosclerosis. Atherosclerosis is a disease that affects arteries. There is a chronic inflammatory reaction in the walls of the arteries with deposition of cholesterol and fatty proteins. This may in turn lead to secondary calcification, with reduction in the diameter of the vessels impeding distal flow. The plaque itself may be a site for attraction of platelets that may fall off embolized distally. Plaque fissuring may occur, which allows fresh clots to form and occlude the vessel. The importance of atherosclerosis and its effects depend upon which vessel is affected. If atherosclerosis occurs in the carotid artery, small emboli may form and produce a stroke. In the heart, plaque fissuring may produce an acute vessel thrombosis, producing a myocardial infarction heart attack. In the legs, chronic narrowing of vessels may limit the ability of the patient to walk and ultimately cause distal ischemia and gangrene of the toes. In the clinic, varicose veins. Varicose veins are tortuous dilated veins that typically occur in the legs, although they may occur in the superficial veins of the arm and in other organs. In normal individuals, the movement of adjacent leg muscles pumps the blood in the veins to the heart. Blood is also pumped from the superficial veins through the investing layer of fascia of the leg into the deep veins. Valves in these perforating veins may become damaged, allowing blood to pass in the opposite direction. This increased volume and pressure produces dilatation and tortuosity of the superficial veins, figure 1.27. Apart from the unsightliness of larger veins, the skin may become pigmented and atrophic with a poor response to tissue trauma. In some patients, even small trauma may produce skin ulceration, which requires elevation of the limb and application of pressure bandages to heal. Treatment of varicose veins depends on their location, size, and severity. Typically, the superficial varicose veins can be excised and stripped, allowing blood only to drain into the deep system. Varicose veins. Figure 1.27 photograph demonstrating varicose veins. In the clinic, anastomosis and collateral circulation. All organs require a blood supply from the arteries and drainage by veins. Within most organs, there are multiple ways of perfusing the tissue such that if the main vessel feeding the organ or vein draining the organ is blocked, a series of smaller vessels, collateral vessels, continue to supply and drain the organ. In certain circumstances, organs have more than one vessel perfusing them, such as the hand, which is supplied by the radial and ulnar arteries. Loss of either the radial or the ulnar artery may not produce any symptoms of reduced perfusion to the hand. There are circumstances in which loss of a vein produces significant venous collateralization. Some of these venous collaterals become susceptible to bleeding. This is a considerable problem in patients who have undergone portal vein thrombosis or occlusion, where venous drainage from the gut bypasses the liver through collateral veins to return to the systemic circulation. Normal vascular anastomosis associated with an organ are important. Some organs, such as the duodenum, have a dual blood supply arising from the branches of the celiac trunk and also from the branches of the superior mesenteric artery. Should either of these vessels be damaged, blood supply will be maintained to the organ. The brain has multiple vessels supplying it, dominated by the carotid arteries and the vertebral arteries. Vessels within the brain are end arteries and have a poor collateral circulation, hence any occlusion will produce long-term cerebral damage. Lymphatic system, lymphatic vessels. Lymphatic vessels form an extensive and complex interconnected network of channels which begin as porous blind-ended lymphatic capillaries in tissues of the body and converge to form a number of larger vessels, which ultimately connect with large veins in the root of the neck. Lymphatic vessels mainly collect fluid lost from vascular capillary beds during nutrient exchange processes and deliver it back to the venous side of the vascular system, figure 1.28. Also included in this interstitial fluid that drains into the lymphatic capillaries are pathogens, cells of the lymphocytic system, cell products such as hormones, and cell debris. In the small intestine, certain fats absorbed and processed by the intestinal epithelium are packaged into protein-coated lipid droplets, chylomicrons, which are released from the epithelial cells and enter the interstitial compartment. Together with other components of the interstitial fluid, the chylomicrons drain into lymphatic capillaries known as lacteals in the small intestine and are ultimately delivered to the venous system in the neck. The lymphatic system is therefore also a major route of transport for fat absorbed by the gut. The fluid in most lymphatic vessels is clear and colorless and is known as lymph. That carried by lymphatic vessels from the small intestine is opaque and milky because of the presence of chylomicrons and is termed chyle. There are lymphatic vessels in most areas of the body, including those associated with the central nervous system, Louvo A. al. Nature 2015, 523, 337-41, Aspelund A. et al., JXP Med 2015, 212, 991-9. Exceptions include bone marrow and avascular tissue such as epithelia and cartilage. The movement of lymph through the lymphatic vessels is generated mainly by the indirect action of adjacent structures, particularly by contraction of skeletal muscles and pulses in arteries. Unidirectional flow is maintained by the presence of valves in the vessels. Figure 1.28. Lymphatic vessels mainly collect fluid lost from vascular capillary beds during nutrient exchange processes and deliver it back to the venous side of the vascular system, lymph nodes. Lymph nodes are small, 0.1 to 2.5 cm long, encapsulated structures that interrupt the course of lymphatic vessels and contain elements of the body's defense system, such as clusters of lymphocytes and macrophages. They act as elaborate filters that trap and phagocytose particulate matter in the lymph that percolates through them. In addition, they detect and defend against foreign antigens that are also carried in the lymph. Figure 1.28. Because lymph nodes are efficient filters and flow through them is slow, cells that metastasize migrate away from primary tumors and enter lymphatic vessels often lodge and grow as secondary tumors in lymph nodes. Lymph nodes that drain regions that are infected or contain other forms of disease can enlarge or undergo certain physical changes, such as becoming hard or tender. These changes can be used by clinicians to detect pathologic changes or to track spread of disease. A number of regions in the body are associated with clusters or particular abundance of lymph nodes. Figure 1.29. Not surprisingly, nodes in many of these regions drain the body's surface, the digestive system, or the respiratory system. All three of these areas are high-risk sites for the entry of foreign pathogens. Lymph nodes are abundant and accessible to palpation in the axilla, the groin and femoral region, and the neck. Deep sites that are not palpable include those associated with the trachea and bronchi in the thorax, and with the aorta and its branches in the abdomen. Lymphatic trunks and ducts. All lymphatic vessels coalesce to form larger trunks or ducts, which drain into the venous system at sites in the neck where the internal jugular veins join the subclavian veins to form the brachiocephalic veins. Figure 1.30. Lymph from the right side of the head and neck, the right upper limb, and the right side of the thorax is carried by lymphatic vessels that connect with veins on the right side of the neck. Lymph from all other regions of the body is carried by lymphatic vessels that drain into veins on the left side of the neck. Specific information about the organization of the lymphatic system in each region of the body is discussed in the appropriate chapter. Figure 1.2. 9 regions associated with clusters or a particular abundance of lymph nodes. The neck. In the clinic, lymph nodes. Lymph nodes are efficient filters and have an internal honeycomb of reticular connective tissue filled with lymphocytes. These lymphocytes act on bacteria, viruses, and other bodily cells to destroy them. Lymph nodes tend to drain specific areas, and if infection occurs within a drainage area, the lymph node will become active. The rapid cell turnover and production of local inflammatory mediators may cause the node to enlarge and become tender. Similarly, in patients with malignancy, the lymphatics may drain metastasizing cells to the lymph nodes. These can become enlarged and inflamed and will need to be removed if clinically symptomatic. Lymph nodes may become diffusely enlarged in certain systemic illnesses, e.g., viral infection, or local groups may become enlarged with primary lymph node malignancies, such as lymphoma. Figure 1.31. figure 1.31a. This computed tomogram with contrast in the axial plane demonstrates the normal, common carotid arteries and internal jugular veins with numerous other non-enhancing nodules that represent lymph nodes in a patient with lymphoma. B. This computed tomogram with contrast in the axial plane demonstrates a large anterior soft tissue mediastinal mass that represents a lymphoma. Nervous system. The nervous system can be separated into parts based on structure and on function. Structurally, it can be divided into the central nervous system, CNS, and the peripheral nervous system, PNS, figure 1.32 system. Functionally, it can be divided into somatic and visceral parts. The CNS is composed of the brain and spinal cord, both of which develop from the neural tube in the embryo. The PNS is composed of all nervous structures outside the CNS that connect the CNS to the body. Elements of this system developed from neural crest cells and as outgrowths of the CNS. The PNS consists of the spinal and cranial nerves, visceral nerves and plexuses, and the enteric system. The detailed anatomy of a typical spinal nerve is described in Chapter 2, as is the way spinal nerves are numbered. Cranial nerves are described in Chapter 8. The details of nerve plexuses are described in chapters dealing with the specific regions in which the plexuses are located. Central nervous system, brain. The parts of the brain are the cerebral hemispheres, the cerebellum, and the brainstem. The cerebral hemispheres, the body, figure 1.32 CNS and PNS, consist of an outer portion, or the gray matter, containing cell bodies, and inner portion, or the white matter, made up of axons forming tracks or pathways, and the ventricles, which are spaces filled with CSF. The cerebellum has two lateral lobes and a midline portion. The components of the brainstem are classically defined as the diencephalon, midbrain, pons, and medulla. However, in common usage today, the term brainstem usually refers to the midbrain, pons, and medulla. A further discussion of the brain can be found in Chapter 8, Spinal cord. The spinal cord is the part of the CNS in the superior two-thirds of the vertebral canal. It is roughly cylindrical in shape and is circular to oval in cross-section with a central canal. A further discussion of the spinal cord can be found in Chapter 2. Meninges. The meninges, figure 1.33, are three connective tissue coverings that surround, protect, and suspend the brain and spinal cord within the cranial cavity and vertebral canal, respectively. The dura mater is the thickest and most external of the coverings. The arachnoid matter is against the internal surface of the dura mater, and the pia mater is adherent to the brain and spinal cord. Between the arachnoid and pia mater is the subarachnoid space, which contains CSF. A further discussion of the cranial meninges can be found in Chapter 8, and of the spinal meninges in Chapter 2, functional subdivisions of the CNS. Functionally, the nervous system can be divided into somatic and visceral parts. Figure 1.3, arrangement of meninges in the cranial cavity. The somatic part. Soma, from the Greek for body, innervate structures, skin, and most skeletal muscle, derived from somites in the embryo, and is mainly involved with receiving and responding to information from the external environment. The visceral part. Viscera, from the Greek for guts, innervates organ systems in the body and other visceral elements such as smooth muscle and glands in peripheral regions of the body. It is concerned mainly with detecting and responding to information from the internal environment. Somatic part of the nervous system. The somatic part of the nervous system consists of nerves that carry conscious sensations from peripheral regions back to the CNS, and in nerves that innervate voluntary muscles. Somatic nerves arise segmentally along the developing CNS in association with somites, which are themselves arranged segmentally along each side of the neural tube, figure 1.34. Part of each somite, the dermatomyotome, gives rise to skeletal muscle and the dermis of the skin. As cells of the dermatomyotome differentiate, they migrate into posterior, dorsal, and anterior ventral areas of the developing body. Cells that migrate anteriorly give rise to muscles of the limbs and trunk, hypaxial muscles, and to the associated dermis. And cells that migrate posteriorly give rise to the intrinsic muscles of the back, apaxial muscles, and the associated dermis. Developing nerve cells within anterior regions of the neural tube extend processes peripherally into posterior and anterior regions of the differentiating dermatomyotome of each somite. Simultaneously, derivatives of neural crest cells derived from neural folds during formation of the neural tube differentiate into neurons on each side of the neural tube and extend processes both medially and laterally. Figure 1.35. Medial processes pass into the posterior aspect of the neural tube, and lateral processes pass into the differentiating regions of the adjacent dermatomyotome. Neurons that develop from cells within the spinal cord are motor neurons, and those that develop from neural crest cells are sensory neurons. Somatic sensory and somatic motor fibers that are organized segmentally along the neural tube become parts of all spinal nerves and some cranial nerves. The clusters of sensory nerve cell bodies derived from neural crest cells and located outside the CNS form sensory ganglia. Generally, all sensory information passes into the posterior aspect of the spinal cord, and all motor fibers leave anteriorly. Somatic sensory neurons carry information from the periphery into the CNS and are also called somatic sensory afferents or general somatic afferents, GSAs. The modalities carried by these nerves include temperature, pain, touch, and proprioception. Proprioception is the sense of determining the position and movement of the musculoskeletal system detected by special receptors in muscles and tendons. Somatic motor fibers carry information away from the CNS to skeletal muscles and are also called somatic motor efferents or general somatic efferents, GSEs. Like somatic sensory fibers that come from the periphery, somatic motor fibers can be very long. They extend from cell bodies in the spinal cord to the muscle cells they innervate, dermatomes. Because cells from a specific somite develop into the dermis of the skin in a precise location, somatic sensory fibers originally associated with that somite enter the posterior. Figure 1.35, somatic sensory and motor neurons. Blue lines indicate motor nerves and red lines indicate sensory nerves. 32. Region of the spinal cord at a specific level and become part of one specific spinal nerve. Figure 1.36. Each spinal nerve therefore carries somatic sensory information from a specific area of skin on the surface of the body. A dermatome is that area of skin supplied by a single spinal cord level or on one side by a single spinal nerve. There is overlap in the distribution of dermatomes, but usually a specific region within each dermatome can be identified as an area supplied by a single spinal cord level. Testing touch in these autonomous zones in a conscious patient can be used to localize lesions to a specific spinal nerve or to a specific level in the spinal cord. Myotomes, somatic motor nerves that were originally associated with a specific somite emerge from the interior region of the spinal cord and, together with sensory nerves from the same level, become part of one spinal nerve. Therefore, each spinal nerve carries somatic motor fibers to muscles that originally developed from the related somite. A myotome is that portion of a skeletal muscle innervated by a single spinal cord level or on one side by a single spinal nerve. Myotomes are generally more difficult to test than dermatomes because each skeletal muscle in the body often develops from more than one somite and is therefore innervated by nerves derived from more than one spinal cord level. Figure 1.37. Testing movements at successive joints can help in localizing lesions to specific nerves or to a specific spinal cord level. For example, muscles that move the shoulder joint are innervated mainly by spinal nerves from spinal cord levels C5 and C6. Muscles that move the elbow are innervated mainly by spinal nerves from spinal cord levels C6 and C7. The muscles in the hand are innervated mainly by spinal nerves from spinal cord levels C8 and T1. Visceral part of the nervous system. The visceral part of the nervous system, as in the somatic part, consists of motor and sensory components. Sensory nerves monitor changes in the viscera, and motor nerves mainly innervate smooth muscle, cardiac muscle, and glands. The visceral motor component is commonly referred to as the autonomic division of the PNS and is subdivided into sympathetic and parasympathetic parts, clinic, dermatomes, and myotomes. A knowledge of dermatomes and myotomes is absolutely fundamental to carrying out a neurological examination. A typical dermatome map is shown in Fig 1.38. Clinically, a dermatome is that area of skin supplied by a single spinal nerve or spinal cord level. A myotome is that region of skeletal muscle innervated by a single spinal nerve or spinal cord level. Most individual muscles of the body are innervated by more than one spinal cord level, so the evaluation of myotomes is usually accomplished by testing movements of joints or muscle groups. Like the somatic part of the nervous system, the visceral part is segmentally arranged and develops in a parallel fashion, Figure 1.39. Visceral sensory neurons that arise from neural crest cells send processes medially into the adjacent neural tube and laterally into regions associated with the developing body. These sensory neurons and their processes, referred to as general visceral afferent fibers, GVAs, are associated primarily with chemoreception, mechanoreception, and stretch reception. Visceral motor neurons that arise from cells in lateral regions of the neural tube send processes out of the anterior aspect of the tube. Unlike in the somatic part, these processes, containing general visceral efferent fibers, GVs, synapse with other cells, usually other visceral motor neurons that develop outside the CNS from neural crest cells that migrate away from their original positions close to the developing neural tube. The visceral motor neurons located in the spinal cord are referred to as preganglionic motor neurons, and their axons are called preganglionic fibers. The visceral motor neurons located outside the CNS are referred to as postganglionic motor neurons, and their axons are called postganglionic fibers. The cell bodies of the visceral motor neurons outside the CNS often associate with each other in a discrete mass called a ganglion. Visceral sensory and motor fibers enter and leave the CNS with their somatic equivalents, Figure 1.40. Visceral sensory fibers enter the spinal cord together with somatic sensory fibers through posterior roots of spinal nerves. Preganglionic fibers of visceral motor neurons exit the spinal cord in the anterior roots of spinal nerves, along with fibers from somatic motor neurons. Postganglionic fibers traveling to visceral elements in the periphery are found in the posterior and anterior rami branches of spinal nerves. Visceral motor and sensory fibers that travel to and from viscera form named visceral branches that are separate from the somatic branches. These nerves generally form plexuses from which arise branches to the viscera. Visceral motor and sensory fibers do not enter and leave the CNS at all levels, Figure 1.41. In the cranial region, visceral components are associated with 4 of the 12 cranial nerves, CN2, 7, IX, and X. In the spinal cord, visceral components are associated mainly with spinal cord levels T1 to L2 and S2 to S4. Visceral motor components associated with spinal levels T1 to L2 are termed sympathetic. Those visceral motor components in cranial and sacral regions on either side of the sympathetic region are termed parasympathetic. The sympathetic system innervates structures in peripheral regions of the body and viscera. The parasympathetic system is more restricted to innervation of the viscera only. Terminology: spinal sympathetic and spinal parasympathetic neurons share certain developmental and phenotypic features that are different from those of cranial parasympathetic neurons. Based on this, some researchers have suggested reclassifying all spinal visceral motor neurons as sympathetic. Espinoza Medina Thurston, Other Science, 2016, 354, 893,897. Others are against reclassification, arguing that the results only indicate that the neurons are spinal in origin. Figure 1.4. One parts of the CNS associated with visceral motor components. Neuhuber W. and others, Anat Rec. 2017, 369 to 1370. In addition, sacral nerves do not enter the sympathetic trunk, nor do they have postganglionic fibers that travel to the periphery on spinal nerves, as do T1L2 visceral motor fibers. We have chosen to retain the classification of S2, 3, 4 visceral motor neurons as parasympathetic. Parasympathetic simply means on either side of the sympathetic, which correctly describes their anatomy. Sympathetic system. The sympathetic part of the autonomic division of the PNS leaves thoracolumbar regions of the spinal cord with the somatic components of spinal nerves T1 to L2, figure 1.42. On each side, a paravertebral sympathetic trunk extends from the base of the skull to the inferior end of the vertebral column, where the two trunks converge anteriorly to the coccyx at the ganglion impar. Each trunk is attached to the anterior rami of spinal nerves and becomes the route by which sympathetics are distributed to the periphery and all viscera. Visceral motor preganglionic fibers leave the T1 to L2 part of the spinal cord in anterior roots. The fibers then enter the spinal nerves, pass through the anterior rami and into the sympathetic trunks. One trunk is located on each side of the vertebral column, paravertebral, and positioned anterior to the anterior rami. Along the trunk is a series of segmentally arranged ganglia, formed from collections of postganglionic neuronal cell bodies, where the preganglionic neurons synapse with postganglionic neurons. Anterior rami of T1 to L2 are connected to the sympathetic trunk or to a ganglion by a white ramus communicans, which carries preganglionic sympathetic fibers and appears white because the fibers it contains are myelinated. Preganglionic sympathetic fibers that enter a paravertebral ganglion or the sympathetic trunk through a white. 1. Peripheral sympathetic innervation at the level of origin of the preganglionic fiber. Preganglionic sympathetic fibers may synapse with postganglionic motor neurons in ganglia associated with the sympathetic trunk, after which postganglionic fibers enter the same anterior ramus and are distributed with peripheral branches of the posterior and anterior rami of that spinal nerve, figure 1.43. The fibers innervate structures at the periphery of the body in regions supplied by the spinal nerve. The gray ramus communicans connects the sympathetic trunk or ganglion to the anterior ramus and contains the postganglionic sympathetic fibers. It appears gray because postganglionic fibers are non-myelinated. The gray ramus communicans is positioned medial to the white ramus communicans. Ramus communicans may take the following 4 pathways to target tissues. Figure 1.4. 4 course of sympathetic nerves that travel to the periphery and spinal nerves that are not the ones through which they left the spinal cord. 2. Peripheral sympathetic innervation above or below the level of origin of the preganglionic fiber. Preganglionic sympathetic fibers may ascend or descend to other vertebral levels where they synapse in ganglia associated with spinal nerves that may or may not have visceral motor input directly from the spinal cord, i.e. those nerves other than T1 to L2, figure 1.44. The postganglionic fibers leave the distant ganglia via gray rami communicantes and are distributed along the posterior and anterior rami of the spinal nerves. The ascending and descending fibers, together with all the ganglia, form the paravertebral sympathetic trunk, which extends the entire length of the vertebral column. The formation of this trunk on each side enables visceral motor fibers of the sympathetic part of the autonomic. Division of the PNS, which ultimately emerge from only a small region of the spinal cord, and 1 to L2 to be distributed to peripheral regions innervated by all spinal nerves. White Rami communicantes only occur in association with spinal nerves T1 to L2, whereas gray Rami communicantes are associated with all spinal nerves. Fibers from spinal cord levels T1 to T5 pass predominantly superiorly, whereas fibers from T5 to L2 pass inferiorly. All sympathetics passing into the head have preganglionic fibers that emerge from spinal cord level T1 and ascend in the sympathetic trunks to the highest ganglion in the neck, the superior cervical ganglion, where they synapse. Postganglionic fibers then travel along blood vessels to target tissues in the head, including blood vessels, sweat glands, small smooth muscles associated with the upper eyelids, and the dilator of the pupil. 3. Sympathetic innervation of thoracic and cervical viscera. Preganglionic sympathetic fibers may synapse with postganglionic motor neurons in ganglia, and then leave the ganglia immediately to innervate thoracic or cervical viscera, figure 1.45. They may ascend in the trunk before synapsing, and after synapsing, the postganglionic fibers may combine with those from other levels to form named visceral nerves, such as cardiac nerves. Often these nerves join branches from the parasympathetic system to form plexuses on or near the surface of the target organ, for example, the cardiac and pulmonary plexuses. Branches of the plexus innervate the organ. Spinal cord levels T1 to T5 mainly innervate cranial, cervical, and thoracic viscera. 4. Sympathetic innervation of the abdomen and pelvic regions and the adrenals. Preganglionic sympathetic fibers may pass through the sympathetic trunk and paravertebral ganglia without synapsing, and together with similar fibers from other levels, form splanchnic nerves greater, lesser, least, lumbar, and sacral, which pass into the abdomen and pelvic regions, figure 1.46. The preganglionic fibers in these nerves are derived from spinal cord levels T5 to L2. The splanchnic nerves generally connect with sympathetic ganglia around the roots of major arteries that branch from the abdominal aorta. These ganglia are part of a large prevertebral plexus that also has input from the parasympathetic part of the autonomic division of the PNS. Postganglionic sympathetic fibers are distributed in extensions of this plexus, predominantly along arteries, to viscera in the abdomen and pelvis. Some of the preganglionic fibers in the prevertebral plexus do not synapse in the sympathetic ganglia of the plexus, but pass through the system to the adrenal gland, where they synapse directly with cells of the adrenal medulla. These cells are homologs of sympathetic postganglionic neurons and secrete adrenaline and noradrenaline into the vascular system, parasympathetic system, the parasympathetic part of the autonomic division of the PNS, figure 1.47, leaves cranial and sacral regions of the CNS in association with figure 1.47, parasympathetic part of the autonomic division of the PNS. The body and cranial nerves 2, 7, IX and X2, 7 and IX carry parasympathetic fibers to structures within the head and neck only, whereas X, the vagus nerve, also innervates thoracic and most abdominal viscera, and in spinal nerves S2 to S4, sacral parasympathetic fibers innervate inferior abdominal viscera, pelvic viscera, and the arteries associated with erectile tissues of the perineum. Like the visceral motor nerves of the sympathetic part, the visceral motor nerves of the parasympathetic part generally have 2 neurons in the pathway. The preganglionic neurons are in the CNS, and fibers leave in the cranial nerves, sacral preganglionic parasympathetic fibers. In the sacral region, the preganglionic parasympathetic fibers form special visceral nerves, the pelvic splanchnic nerves, which originate from the anterior rami of S2 to S4, and interpelvic extensions of the large prevertebral plexus formed around the abdominal aorta. These fibers are distributed to pelvic and abdominal viscera, mainly along blood vessels. The postganglionic motor neurons are in the walls of the viscera. In organs of the gastrointestinal system, preganglionic fibers do not have a postganglionic parasympathetic motor neuron in the pathway. Instead, preganglionic fibers synapse directly on neurons in the ganglia of the enteric system. Cranial nerve, preganglionic parasympathetic fibers. The preganglionic parasympathetic motor fibers in CN2, 7, and IX separate from the nerves and connect with one of 4 distinct ganglia, which house postganglionic motor neurons. These 4 ganglia are near major branches of CN5 postganglionic fibers, leave the ganglia, join the branches of CNV, and are carried to target tissues, salivary, mucous, and lacrimal glands, constrictor muscle of the pupil, and ciliary muscle in the eye. With these branches, the vagus nerve X gives rise to visceral branches along its course. These branches contribute to plexuses associated with thoracic viscera or to the large prevertebral plexus in the abdomen and pelvis. Many of these plexuses also contain sympathetic fibers. When present, postganglionic parasympathetic neurons are in the walls of the target viscera. Visceral sensory innervation, visceral afferents. Visceral sensory fibers generally accompany visceral motor fibers. Visceral sensory fibers accompany sympathetic fibers. Visceral sensory fibers follow the course of sympathetic fibers entering the spinal cord at similar spinal cord levels. However, visceral sensory fibers may also enter the spinal cord at levels other than those associated with motor output. For example, visceral sensory fibers from the heart may enter at levels higher than spinal cord level T1. Visceral sensory fibers that accompany sympathetic fibers are mainly concerned with detecting pain. Visceral sensory fibers accompany parasympathetic fibers. Visceral sensory fibers accompanying parasympathetic fibers are carried mainly in IX and X and in spinal nerves S2 to S4. Visceral sensory fibers in IX carry information from chemoreceptors and baroreceptors associated with the walls of major arteries in the neck and from receptors in the pharynx. Visceral sensory fibers in X include those from cervical viscera and major vessels and viscera in the thorax and abdomen. Visceral sensory fibers from pelvic viscera and the distal parts of the colon are carried in S2 to S4. Visceral sensory fibers associated with parasympathetic fibers primarily relay information to the CNS about the status of normal physiological processes and reflex activities. The enteric system. The enteric nervous system consists of motor and sensory neurons and their support cells, which form 2 interconnected plexuses, the myenteric and submucous nerve plexuses. Within the walls of the gastrointestinal tract, figure 1.48, each of these plexuses is formed by ganglia, which house the nerve cell bodies and associated cells, and bundles of nerve fibers which pass between ganglia and from the ganglia into surrounding tissues. Neurons in the enteric system are derived from neural crest cells originally associated with occipitocervical and sacral regions. Interestingly, more neurons are reported to be in the enteric system than in the spinal cord itself. Sensory and motor neurons within the enteric system control reflex activity within and between parts of the gastrointestinal system. These reflexes regulate peristalsis, secretomotor activity, and vascular tone. These activities can occur independently of the brain and spinal cord, but can also be modified by input from preganglionic, parasympathetic, and postganglionic sympathetic fibers. Sensory information from the enteric system is carried back to the CNS by visceral sensory fibers. Nerve plexuses. Nerve plexuses are either somatic or visceral and combine fibers from different sources or levels to form new nerves with specific targets or destinations. Figure 1.49. Plexuses of the enteric system also generate reflex activity independent of the CNS. Somatic plexuses. Major somatic plexuses formed from the anterior ramiospinal nerves are the cervical C1 to C4, brachial C5 to T1, lumbar L1 to L4, sacral L4 to S4, and coccygeals 5 to co plexuses. Except for spinal nerve T1, The anterior rami of thoracic spinal nerves remain independent and do not participate in plexuses. Visceral plexuses. Visceral nerve plexuses are formed in association with viscera and generally contain efferent sympathetic and parasympathetic and afferent components, figure 1.49. These plexuses include cardiac and pulmonary plexuses in the thorax and a large prevertebral plexus in the abdomen anterior to the aorta, which extends inferiorly onto the lateral walls of the pelvis. The massive prevertebral plexus supplies input to and receives output from all abdominal and pelvic viscera. In the clinic, referred pain occurs when sensory information comes to the spinal cord from one location, but is interpreted by the CNS as coming from another location innervated by the same spinal cord level. Usually this happens when the pain information comes from a region, such as the gut, which has a low amount of sensory output. These afferents converge on neurons at the same spinal cord level that receive information from the skin, which is an area with a high amount of sensory output. As a result, pain from the normally low output region is interpreted as coming from the normally high output region. Pain is most often referred from a region innervated by the visceral part of the nervous system to a region innervated at the same spinal cord level by the somatic side of the nervous system. Pain can also be referred from one somatic region to another. For example, irritation of the peritoneum on the inferior surface of the diaphragm, which is innervated by the phrenic nerve, can be referred to the skin on the top of the shoulder, which is innervated by other somatic nerves arising at the same spinal cord level. Other systems. Specific information about the organization and components of the respiratory, gastrointestinal, and urogenital systems will be discussed in each of the succeeding chapters of this text. Somatic plexuses, clinical cases. Case 1, appendicitis. A young man sought medical care because of central abdominal pain that was diffuse and colicky. After some hours, the pain began to localize in the right iliac fossa and became constant. He was referred to an abdominal surgeon who removed a grossly inflamed appendix. The patient made an uneventful recovery. When the appendix becomes inflamed, the visceral sensory fibers are stimulated. These fibers enter the spinal cord with the sympathetic fibers at spinal cord level T10. The pain is referred to the dermatome of T10, which is in the umbilical region, figure 1.50. The pain is diffuse, not focal. Every time a peristaltic wave passes through the ileocecal region, the pain recurs. This intermittent type of pain is referred to as colic. In the later stages of the disease, the appendix contacts and irritates the parietal peritoneum and the right iliac fossa, which is innervated by somatic sensory nerves. This produces a constant focal pain, which predominates over the colicky pain that the patient felt some hours previously. The patient no longer interprets the referred pain from the T10 dermatome. Although this is a typical history for appendicitis, it should always be borne in mind that the patient's symptoms and signs may vary. The appendix is situated in a retrocecal position in approximately 70% of patients. Therefore, it may never contact the parietal peritoneum anteriorly in the right iliac fossa. It is also possible that the appendix is long and may directly contact other structures. As a consequence, the patient may have other symptoms, e.g., the appendix may contact the ureter, and the patient may then develop urological symptoms. Although appendicitis is common, other disorders, for example of the bowel and pelvis, may produce similar symptoms. Figure 1.50 mechanism for referred pain from an inflamed appendix to the T10 dermatome. Conceptual overview. General description. The back consists of the posterior aspect of the body and provides the musculoskeletal axis of support for the trunk. Bony elements consist mainly of the vertebrae, although proximal elements of the ribs, superior aspects of the pelvic bones, and posterior basal regions of the skull contribute to the back skeletal framework, figure 2.1. Associated muscles interconnect the vertebrae and ribs with each other and with the pelvis and skull. The back contains the spinal cord and proximal parts of the spinal nerves, which send and receive information to and from most of the body. Functions. Support. Skeletal and muscular elements of the back support the body's weight transmit forces through the pelvis to the lower limbs, carry and position the head, and brace and help maneuver the upper limbs. The vertebral column is positioned posteriorly in the body at the midline. When viewed laterally, it has a number of curvatures, figure 2.2. The primary curvature of the vertebral column is concave anteriorly, reflecting the original shape of the embryo, and is retained in the thoracic and sacral regions in adults. And secondary curvatures, which are concave posteriorly, form in the cervical and lumbar regions and bring the center of gravity into a vertical line, which allows the body's weight to be balanced on the vertebral column in a way that expends the least amount of muscular energy to maintain an upright bipedal stance. As stresses on the back increase from the cervical to lumbar regions, lower back problems are common. Movement. Muscles of the back consist of extrinsic and intrinsic groups. The extrinsic muscles of the back move the upper limbs and the ribs. The intrinsic muscles of the back maintain posture and move the vertebral column. These movements include flexion, anterior bending, extension, lateral flexion, and rotation, figure 2.3. Although the amount of movement between any two vertebrae is limited, the effects between vertebrae are additive along the length of the vertebral column. Also, freedom of movement and extension are limited in the thoracic region relative to the lumbar part of the vertebral column. Muscles in more anterior regions flex the vertebral column, early embryo. In the cervical region, the first two vertebrae and associated muscles are specifically modified to support and position the head. The head flexes and extends in the nodding motion on vertebra CI, and rotation of the head occurs as vertebra CI moves on vertebra C, figure 2.3. Protection of the nervous system. The vertebral column and associated soft tissues of the back contain the spinal cord and proximal parts of the spinal nerves, figure 2.4. The more distal parts of the spinal nerves pass into all other regions of the body, including certain regions of the head. Component parts. Bones. The major bones of the back are the 33 vertebrae, figure 2.5. The number and specific characteristics of the vertebrae vary depending on the body region with which they are associated. There are 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 3 to 4 coccygeal vertebrae. The sacral vertebrae fuse into a single bony element, the sacrum. The coccygeal vertebrae are rudimentary in structure, vary in number from 3 to 4, and often fuse into a single coccyx. Typical vertebra. A typical vertebra consists of a vertebral body and a vertebral arch, figure 2.6. The vertebral body is anterior and is the major weight-bearing component of the bone. It increases in size from vertebra CII to vertebra LV. Fibrocartilaginous intervertebral discs separate the vertebral bodies of adjacent vertebrae. The vertebral arch is firmly anchored to the posterior surface of the vertebral body by 2 pedicles, which form the lateral pillars of the vertebral arch. The roof of the vertebral arch is formed by right and left laminae, which fuse at the midline. The vertebral arches of the vertebrae are aligned to form the lateral and posterior walls of the vertebral canal, which extends from the first cervical vertebra CI to the last sacral vertebra SV. This bony canal contains the spinal cord and its protective membranes, together with blood vessels, connective tissue, fat, and proximal parts of spinal nerves. The vertebral arch of a typical vertebra has a number of characteristic projections which serve as attachments for muscles and ligaments, and levers for the action of muscles, and sites of articulation with adjacent vertebrae. A spinous process projects posteriorly and generally inferiorly from the roof of the vertebral arch. On each side of the vertebral arch, a transverse process extends laterally from the region where a lamina meets a pedicle. From the same region, a superior articular process and an inferior articular process articulate with similar processes on adjacent vertebrae. Each vertebra also contains rib elements. In the thorax, these costal elements are large and form ribs, which articulate with the vertebral bodies and transverse processes. In all other regions, these rib elements are small and are incorporated into the transverse processes. Occasionally, they develop into ribs in regions other than the thorax, usually in the lower cervical and upper lumbar regions. Muscles. Muscles in the back can be classified as extrinsic or intrinsic based on their embryological origin and type of innervation, figure 2.7. The extrinsic muscles are involved with movements of the upper limbs and thoracic wall and, in general, are innervated by anterior rami of spinal nerves. The superficial group of these muscles is related to the upper limbs, while the intermediate layer of muscles is associated with the thoracic wall. All of the intrinsic muscles of the back are deep in position and are innervated by the posterior rami of spinal nerves. They support and move the vertebral column and participate in moving the head. One group of intrinsic muscles also moves the ribs relative to the vertebral column, figure 2.6. A typical vertebra, A, superior view, B, lateral view, figure 2.7, back muscles, A, extrinsic muscles, B, intrinsic muscles, vertebral canal. The spinal cord lies within a bony canal formed by adjacent vertebrae and soft tissue elements, the vertebral canal, figure 2.8. The anterior wall is formed by the vertebral bodies of the vertebrae, intervertebral discs, and associated ligaments. The lateral walls and roof are formed by the vertebral arches and ligaments. Within the vertebral canal, the spinal cord is surrounded by a series of 3 connective tissue membranes, the meninges, and the pia mater is the innermost membrane and is intimately associated with the surface of the spinal cord. On the second membrane, the arachnoid mater is separated from the pia by the subarachnoid space, which contains cerebrospinal fluid. In the thickest and most external of the membranes, the dura mater lies directly against, but is not attached to, the arachnoid mater. In the vertebral canal, the dura mater is separated from surrounding bone by an extradural epidural space containing loose connective tissue, fat, and a venous plexus, spinal nerves. The 31 pairs of spinal nerves are segmental in distribution and emerge from the vertebral canal between the pedicles of adjacent vertebrae. There are 8 pairs of cervical nerves C1 to C8, 12 thoracic 1 to T12, 5 lumbar L1 to L5, 5 sacrals 1 to S5, and 1 coccygeal co. Each nerve is attached to the spinal cord by a posterior root and an anterior root, figure 2.9. After exiting the vertebral canal, each spinal nerve branches into a posterior ramus. Collectively, the small posterior rami innervate the back end, and anterior ramus. The much larger anterior rami innervate most other regions of the body except the head, which is innervated predominantly but not exclusively by cranial nerves. The anterior rami form the major somatic plexuses, cervical, brachial, lumbar, and sacral of the body. Major visceral components of the PNS sympathetic trunk and prevertebral plexus of the body are also associated mainly with the anterior rami of spinal nerves. Relationship to other regions. Head, cervical regions of the back constitute the skeletal and much of the muscular framework of the neck, which in turn supports and moves the head, figure 2.10. The brain and cranial meninges are continuous with the spinal cord meninges at the foramen magnum of the skull. The paired vertebral arteries ascend, one on each side, through foramina in the transverse processes of cervical vertebrae, and pass through the foramen magnum to participate with the internal carotid arteries in supplying blood to the brain, thorax, abdomen, and pelvis. The different regions of the vertebral column contribute to the skeletal framework of the thorax, abdomen, and pelvis, figure 2.1. In addition to providing support for each of these parts of the body, the vertebrae provide attachments for muscles and fascia and articulation sites for other bones. The anterior rami of spinal nerves associated with the thorax, abdomen, and pelvis pass into these parts of the body from the back. Limbs. The bones of the back provide extensive attachments for muscles associated with anchoring and moving the upper limbs on the trunk. This is less true of the lower limbs, which are firmly anchored to the vertebral column through articulation of the pelvic bones with the sacrum. The upper and lower limbs are innervated by anterior rami of spinal nerves that emerge from cervical and lumbosacral levels, respectively, of the vertebral column. Key features: long vertebral column and short spinal cord. During development, the vertebral column grows much faster than the spinal cord. As a result, the spinal cord does not extend the entire length of the vertebral canal, figure 2.1. In the adult, the spinal cord typically ends between vertebrae lee and lei, although it can end as high as vertebrae txii and as low as the disc between vertebrae lee and lee. Spinal nerves originate from the spinal cord at increasingly oblique angles from vertebrae ci to co, and the nerve roots pass in the vertebral canal for increasingly longer distances. Their spinal cord level of origin therefore becomes increasingly dissociated from their vertebral column level of exit. This is particularly evident for lumbar and sacral spinal nerves. Figure 2.1. One vertebral canal, spinal cord, and spinal nerves. Intervertebral foramina and spinal nerves. Each spinal nerve exits the vertebral canal laterally through an intervertebral foramen, figure 2.12. The foramen is formed between adjacent vertebral arches and is closely related to intervertebral joints. The superior and inferior margins are formed by notches in adjacent pedicles, and the posterior margin is formed by the articular processes of the vertebral arches and the associated joint. And the anterior border is formed by the intervertebral disc between the vertebral bodies of the adjacent vertebrae. Any pathology that occludes or reduces the size of an intervertebral foramen, such as bone loss, herniation of the intervertebral disc, or dislocation of the zygapophyseal joint, the joint between the articular processes, can affect the function of the associated spinal nerve. Innervation of the back. Posterior branches of spinal nerves innervate the intrinsic muscles of the back and adjacent skin. The cutaneous distribution of these posterior rami extends into the gluteal region of the lower limb and the posterior aspect of the head. Parts of dermatomes innervated by the posterior rami of spinal nerves are shown in figure 2.13. The dorsal rami of L4 and L5 may not have cutaneous branches and may therefore not be represented as dermatomes on the back. Figure 2.1. 3 dermatomes innervated by posterior rami of spinal nerves. Regional anatomy, skeletal framework. Skeletal components of the back consist mainly of the vertebrae and associated intervertebral discs. The skull, scapulae, pelvic bones, and ribs also contribute to the bony framework of the back and provide sites for muscle attachment. Vertebrae, there are approximately 33 vertebrae, which are subdivided into 5 groups based on morphology and location, figure 2.14. The 7 cervical vertebrae between the thorax and skull are characterized mainly by their small size and the presence of a foramen in each transverse process, figs 2.14 and 2.15. 12 thoracic vertebrae are characterized by their articulated ribs, figs 2.14 and 2.16. Although all vertebrae have rib elements, these elements are small and are incorporated into the transverse processes in regions other than the thorax. But in the thorax, the ribs are separate bones and articulate via synovial joints with the vertebral bodies and transverse processes of the associated vertebrae. Inferior to the thoracic vertebrae are 5 lumbar vertebrae, which form the skeletal support for the posterior abdominal wall and are characterized by their large size, figs 2.14 and 2.17. And next are 5 sacral vertebrae fused into one single bone called the sacrum, which articulates on each side with a pelvic bone and is a component of the pelvic wall. Inferior to the sacrum is a variable number, usually 4, of coccygeal vertebrae, which fuse into a single small triangular bone called the coccyx. In the embryo, the vertebrae are formed intersegmentally from cells called sclerotomes, which originate from adjacent somites, figure 2.18. Each vertebra is derived from the cranial parts of the two somites below, one on each side, and the caudal parts of the two somites above. The 64 Fig. 2.16 radiograph of thoracic region of vertebral column. A. Anteroposterior view. B. Lateral view. Figure 2.17 radiograph of lumbar region of vertebral column. A. Anteroposterior view. B. Lateral view. Figure 2.1. A development of the vertebrae. Spinal nerves develop segmentally and pass between the forming vertebrae. Typical vertebra. Typical vertebra consists of a vertebral body and a posterior vertebral arch. Figure 219. Extending from the vertebral arch are a number of processes for muscle attachment and articulation with adjacent bone. The vertebral body is the weight-bearing part of the vertebra and is linked to adjacent vertebral bodies by intervertebral discs and ligaments. The size of vertebral bodies increases inferiorly as the amount of weight supported increases. The vertebral arch forms the lateral and posterior parts of the vertebral foramen. The vertebral foramina of all the vertebrae together form the vertebral canal, which contains and protects the spinal cord. Superiorly, the vertebral canal is continuous through the foramen magnum of the skull, the cranial cavity of the head. The vertebral arch of each vertebra consists of pedicles and laminae. Figure 2.19, and the two pedicles are bony pillars that attach the vertebral arch to the vertebral body. And two laminae are flat sheets of bone that extend from each pedicle to meet in the midline and form the roof of the vertebral arch. A spinous process projects posteriorly and inferiorly from the junction of the two laminae and is a site for muscle and ligament attachment. A transverse process extends posterolaterally from the junction of the pedicle and lamina on each side and is a site for muscle and ligament attachment and for articulation with ribs in the thoracic region, also projecting from the region where the pedicles join the lamina are superior and inferior articular processes, figure 2.19, which articulate with the inferior and superior articular processes respectively of adjacent vertebrae. Between the vertebral body and the origin of the articular processes, each pedicle is notched on its superior and inferior surfaces. These superior and inferior vertebral notches participate in forming intervertebral foramina, cervical vertebrae. The 7 cervical vertebrae are characterized by their small size and by the presence of a foramen in each transverse process. A typical cervical vertebra has the following features. Figure 2.20a. The vertebral body is short in height and square-shaped when viewed from above, and has a concave superior surface and a convex inferior surface. Each transverse process is trough-shaped and perforated by a round foramen transversarium. The spinous process is short and bifid, and the vertebral foramen is triangular. The first and second cervical vertebrae, the atlas and axis, are specialized to accommodate movement of the head. Figure 2.20, continued. Figure 2.20, cond E, sacrum, F coccyx, atlas and axis. Vertebra CI, the atlas articulates with the head. Figure 2.21. Its major distinguishing feature is that it lacks a vertebral body. Figure 2.20b. In fact, the vertebral body of CI fuses onto the body of CII during development to become the dens of CII. As a result, there is no intervertebral disc. Figure 2.21 radiograph showing CI atlas and CI axis vertebrae. Open mouth anteroposterior odontoid peg view between CI and CII. When viewed from above, the atlas is ring-shaped and composed of 2 lateral masses, interconnected by an anterior arch and a posterior arch. Each lateral mass articulates above with an occipital condyle of the skull and below with the superior articular process of vertebra C, the axis. The superior articular surfaces are bean-shaped and concave, whereas the inferior articular surfaces are almost circular and flat. The atlanto-occipital joint allows the head to nod up and down on the vertebral column. The posterior surface of the anterior arch has an articular facet for the dens, which projects superiorly from the vertebral body of the axis. The dens is held in position by a strong transverse ligament of atlas posterior to it, and spanning the distance between the oval attachment facets on the medial surfaces of the lateral masses of the atlas. The dens acts as a pivot that allows the atlas and attached head to rotate on the axis, side to side. Transverse processes of the atlas are large and protrude further laterally than those of the other cervical vertebrae and act as levers for muscle action, particularly for muscles that move the head at the atlantoaxial joints. The axis is characterized by the large tooth-like dens, which extend superiorly from the vertebral body, figs 2.2 billions and 2.2. The anterior surface of the dens has an oval facet for articulation with the anterior arch of the atlas. The two superolateral surfaces of the dens possess circular impressions that serve as attachment sites for strong alar ligaments, one on each side, which connect the dens to the medial surfaces of the occipital condyles. These alar ligaments check excessive rotation of the head and atlas relative to the axis. Thoracic vertebrae articulation with ribs. Typical thoracic vertebra has two partial facets, superior and inferior costal facets on each side of the vertebral body for articulation with the head of its own rib and the head of the rib below, figure 2.20c. The superior costal facet is much larger than the inferior costal facet. The 12 thoracic vertebrae are all characterized by their each transverse process also has a facet transverse costal facet for articulation with the tubercle of its own rib. The vertebral body of the vertebra is somewhat heart-shaped when viewed from above, and the vertebral foramen is circular. Lumbar vertebrae. The 5 lumbar vertebrae are distinguished from vertebrae in other regions by their large size, figure 2.20d. Also, they lack facets for articulation with ribs. The transverse processes are generally thin and long, with the exception of those on vertebra LV, which are massive and somewhat cone-shaped for the attachment of iliolumbar ligaments to connect the transverse processes to the pelvic bones. The vertebral body of a typical lumbar vertebra is cylindrical, and the vertebral foramen is triangular in shape and larger than in the thoracic vertebrae. Sacrum. The sacrum is a single bone that represents the 5 fused sacral vertebrae, figure 2.20e. It is triangular in shape with the apex pointed inferiorly, and is curved so that it has a concave anterior surface and a correspondingly convex posterior surface. It articulates above with vertebra LV and below with the coccyx. It has 2 large L-shaped facets, one on each lateral surface for articulation with the pelvic bones. The posterior surface of the sacrum has 4 pairs of posterior sacral foramina, and the interior surface has 4 pairs of anterior sacral foramina for the passage of the posterior and anterior rami, respectively, of S1 to S4 spinal nerves. The posterior wall of the vertebral canal may be incomplete near the inferior end of the sacrum. Coccyx. The coccyx is a small triangular bone that articulates with the inferior end of the sacrum and represents 3 to 4 fused coccygeal vertebrae, figure 2.20f. It is characterized by its small size and by the absence of vertebral arches and therefore a vertebral canal. Intervertebral foramina. Intervertebral foramina are formed on each side between adjacent parts of vertebrae and associated intervertebral discs, figure 2.2. The foramina allow structures such as spinal nerves and blood vessels to pass in and out of the vertebral canal. An intervertebral foramen is formed by the inferior vertebral notch on the pedicle of the vertebra above and the superior vertebral notch on the pedicle of the vertebra below. The foramen is bordered posteriorly by the zygapophyseal joint between the articular processes of the 2 vertebrae and, figure 2.22, anteriorly by the intervertebral disc and adjacent vertebral bodies. Each intervertebral foramen is a confined space surrounded by bone and ligament and by joints. Pathology in any of these structures and in the surrounding muscles can affect structures within the foramen posterior spaces between vertebral arches. In most regions of the vertebral column, the laminae and spinous processes of adjacent vertebrae overlap to form a reasonably complete bony dorsal wall for the vertebral canal. However, in the lumbar region, large gaps exist between the posterior components of adjacent vertebral arches, figure 2.23. These gaps between adjacent lamina and spinous processes become increasingly wide from vertebra to vertebra LV. The spaces can be widened further by flexion of the vertebral column. These gaps allow relatively easy access to the vertebral canal for clinical procedures. Figure 2.23 spaces between adjacent vertebral arches in the lumbar region in the clinic. Spina bifida. Spina bifida is a disorder in which the two sides of vertebral arches, usually in lower vertebrae, fail to fuse during development, resulting in an open vertebral canal, figure 2.24. There are two types of spina bifida. The commonest type is spina bifida occulta, in which there is a defect in the vertebral arch of LV or psi. This defect occurs in as many as 10% of individuals and results in failure of the posterior arch to fuse in the midline. Clinically, the patient is asymptomatic, although physical examination may reveal a tuft of hair over the spinous processes. A more severe form of spina bifida involves complete failure or fusion of the posterior arch at the lumbosacral junction, with a large outpouching of the meninges. This may contain cerebrospinal fluid, a meningocella, or a portion of the spinal cord, a myelomeningocele. These abnormalities may result in a variety of neurological deficits, including problems with walking and bladder function. Figure 2.24t, one-weighted Mr. image in the sagittal plane demonstrating a lumbosacral myelomeningocele. There is an absence of laminae and spinous processes in the lumbosacral region. In the clinic, vertebroplasty. Vertebroplasty is a relatively new technique in which the body of a vertebra can be filled with bone cement, typically methyl methacrylate. The indications for the technique include vertebral body collapse and pain from the vertebral body, which may be secondary to tumor infiltration. The procedure is most commonly performed for osteoporotic wedge fractures, which are a considerable cause of morbidity and pain in older patients. Osteoporotic wedge fractures, figure 2.25, typically occur in the thoracolumbar region, and the approach to performing vertebroplasty is novel and relatively straightforward. The procedure is performed under sedation or light general. Figure 2.25 radiograph of the lumbar region of the vertebral column, demonstrating a wedge fracture of the L1 vertebra. This condition is typically seen in patients with osteoporosis. Anesthetic. Using X-ray guidance, the pedicle is identified on the anteroposterior image. A metal cannula is placed through the pedicle into the vertebral body. Liquid bone cement is injected via the cannula into the vertebral body, figure 2.26. The function of the bone cement is twofold. First, it increases the strength of the vertebral body and prevents further loss of height. Furthermore, as the bone cement sets, there is a degree of heat generated that is believed to disrupt pain nerve endings. Kyphoplasty is a similar technique that aims to restore some or all of the lost vertebral body height from the wedge fracture by injecting liquid bone cement into the vertebral body. Figure 2.2. 6 radiograph of the lumbar region of the vertebral column, demonstrating 3 intrapedicular needles, all of which have been placed into the middle of the vertebral bodies. The high-density material is radiopaque bone cement, which has been injected as a liquid that will harden. In the clinic, scoliosis. Scoliosis is an abnormal lateral curvature of the vertebral column, figure 2.27. A true scoliosis involves not only the curvature right or left-sided, but also a rotational element of one vertebra upon another. The commonest types of scoliosis are those for which we have little understanding about how or why they occur and are termed idiopathic scoliosis. It is thought that there is some initial axial rotation of the vertebrae, which then alters the locations of the mechanical compressive and distractive forces applied through the vertebral growth plates, leading to changes in speed of bone growth and ultimately changes to spinal curvature. These are never present at birth and tend to occur in either the infantile, juvenile, or adolescent age. Groups. The vertebral bodies and posterior elements, pedicles, and lamina are normal in these patients. When a scoliosis is present from birth, congenital scoliosis, it is usually associated with other developmental abnormalities. In these patients, there is a strong association with other abnormalities of the chest wall, genitourinary tract, and heart disease. This group of patients needs careful evaluation by many specialists. A rare but important group of scoliosis is that in which the muscle is abnormal. Muscular dystrophy is the commonest example. The abnormal muscle does not retain the normal alignment of the vertebral column, and curvature develops as a result. A muscle biopsy is needed to make the diagnosis. Other disorders that can produce scoliosis include bone tumors, spinal cord tumors, and localized disc protrusions. Figure 2.27, severe scoliosis. A. Radiograph, anteroposterior view. B. Volume rendered CT, anterior view, in the clinic. Kyphosis. Kyphosis is abnormal curvature of the vertebral column in the thoracic region, producing a hunchback deformity. This condition occurs in certain disease states, the most dramatic of which is usually secondary to tuberculosis infection of a thoracic vertebral body, where the kyphosis becomes angulated at the site of the lesion. This produces the gibbous deformity, a deformity that was prevalent before the use of antituberculous medication. Figure 2.28, sagittal CT showing kyphosis in the clinic. Lordosis. Lordosis is abnormal curvature of the vertebral column in the lumbar region, producing a swayback deformity in the clinic. Variation in vertebral numbers. There are usually 7 cervical vertebrae, although in certain diseases these may be fused. Fusion of cervical vertebrae. Figure 2.29a can be associated with other abnormalities, for example, Klippel-Feil syndrome, in which there is fusion of vertebrae CI and CII or CV and CVI, and may be associated with a high-riding scapula, Sprengel shoulder, and cardiac abnormalities. Variations in the number of thoracic vertebrae also are well described. One of the commonest abnormalities in the lumbar vertebrae is a partial fusion of vertebra LV with the sacrum, sacralization of the lumbar vertebra. Partial separation of vertebra SI from the sacrum, lumbarization of first sacral vertebra may also occur. Figure 2.29b. The LV vertebra can usually be identified by the iliolumbar ligament, which is a band of connective tissue that runs from the tip of the transverse process of LV to the iliac crest bilaterally. A hemivertebra occurs when a vertebra develops only on one side. Figure 2.29b. Figure 2.2 is vertebral bodies of cervical vertebrae. B. Hemivertebra. C. Axial slice MRI through the LV vertebra. The iliolumbar ligament runs from the tip of the LV vertebra transverse process to the iliac crest in the clinic. The vertebrae and cancer. The vertebrae are common sites for metastatic disease, secondary spread of cancer cells. When cancer cells grow within the vertebral bodies and the posterior elements, they interrupt normal bone cell turnover, leading to either bone destruction or formation, destroying the mechanical properties of the bone. A minor injury may therefore lead to vertebral collapse. Figure 2.30a. Cancer cells have a much higher glucose metabolism compared with normal adjacent bone cells. These metastatic cancer cells can therefore be detected by administering radioisotope-labeled glucose to a patient and then tracing where the labeled glucose has been metabolized. Figure 2.30b. Importantly, vertebrae that contain extensive metastatic disease may extrude fragments of tumor into the vertebral canal, compressing nerves and the spinal cord. Figure 2.30a, MRI of a spine with multiple collapsed vertebrae due to diffuse metastatic myeloma infiltration. B1, B2, positron emission tomography. CT, PET-CT study detecting cancer cells in the spine that have high glucose metabolism in the clinic. Osteoporosis. Osteoporosis is a pathophysiologic condition in which bone quality is normal but the quantity of bone is deficient. It is a metabolic bone disorder that commonly occurs in women in their 50 seconds and 60 seconds and in men in their 70 seconds. Many factors influence the development of osteoporosis, including genetic predetermination, level of activity and nutritional status, and, in particular, estrogen levels in women. Typical complications of osteoporosis include crushed vertebral body fractures, distal fractures of the radius, and hip fractures. Joints between vertebrae in the back. The two major types of joints between vertebrae are and symphysis between vertebral bodies, figure 2.31, and synovial joints between articular processes, figure 2.32. Articular processes. A typical vertebra has a total of 6 joints with adjacent vertebrae, 4 synovial joints, 2 above and 2 below, and 2 symphyses, 1 above and 1 below. Each symphysis includes an intervertebral disc. Although the movement between any 2 vertebrae is limited, the summation of movement among all vertebrae results in a large range of movement by the vertebral column. Movements by the vertebral column include flexion, extension, lateral flexion, rotation, and circumduction. Movements by vertebrae in a specific region, cervical, thoracic, and lumbar, are determined by the shape and orientation of joint surfaces on the articular processes and on the vertebral bodies. With increasing age and poor quality bone, patients are more susceptible to fracture. Healing tends to be impaired in these elderly patients who consequently require long hospital stays and prolonged rehabilitation. Patients likely to develop osteoporosis can be identified by dual photon X-ray absorptiometry DXA scanning. Low-dose X-rays are passed through the bone, and by counting the number of photons detected and knowing the dose given, the number of X-rays absorbed by the bone can be calculated. The amount of X-ray absorption can be directly correlated with the bone mass, and this can be used to predict whether a patient is at risk for osteoporotic fractures. Figure 2.3. 2 zygapophyseal joints, symphyses between vertebral bodies, intervertebral discs. The symphysis between adjacent vertebral bodies is formed by a layer of hyaline cartilage on each vertebral body and an intervertebral disc, which lies between the layers. The intervertebral disc consists of an outer annulus fibrosus, which surrounds a central nucleus pulposus. Figure 2.31. The annulus fibrosus consists of an outer ring of collagen surrounding a wider zone of fibrocartilage arranged in a lamellar configuration. This arrangement of fibers limits rotation between vertebrae. The nucleus pulposus fills the center of the intervertebral disc, is gelatinous, and absorbs compression forces between vertebrae. Degenerative changes in the annulus fibrosus can lead to herniation of the nucleus pulposus. Posterolateral herniation can impinge on the roots of a spinal nerve in the intervertebral foramen, joints between vertebral arches, zygapophyseal joints. The synovial joints between superior and inferior articular processes on adjacent vertebrae are the zygapophyseal joints, figure 2.32. A thin articular capsule attached to the margins of the articular facets encloses each joint. In cervical regions, the zygapophyseal joints slope inferiorly from anterior to posterior, and their shape facilitates flexion and extension. In thoracic regions, the joints are oriented vertically, and their shape limits flexion and extension but facilitates rotation. In lumbar regions, the joint surfaces are curved and adjacent processes interlock, thereby limiting range of movement, though flexion and extension are still major movements in the lumbar region, uncovered vertebral joints. The lateral margins of the upper surfaces of typical cervical vertebrae are elevated into crests or lips termed uncinate processes. These may articulate with the body of the vertebra above to form small uncovertebral synovial joints. Figure 2.3 in the clinic, herniation of intervertebral discs. The discs between the vertebrae are made up of a central portion, the nucleus pulposus, and a complex series of fibrous rings, annulus fibrosus. A tear can occur within the annulus fibrosus, through which the material of the nucleus pulposus can track. After a period of time, this material may track into the vertebral canal or into the intervertebral foramen to impinge on neural structures. In the clinic, back pain. Back pain is an extremely common disorder. It can be related to mechanical problems or to disc protrusion impinging on a nerve. In cases involving discs, it may be necessary to operate and remove the disc that is pressing on the nerve. Not infrequently, patients complain of pain and no immediate cause is found. The pain is therefore attributed to mechanical discomfort, which may be caused by degenerative disease. One of the treatments is to pass a needle into the facet joint and inject it with local anesthetic and corticosteroid. Figure 2.34. This is a common cause of back pain. A disc may protrude posteriorly to directly impinge on the cord or the roots of the lumbar nerves, depending on the level, or may protrude posterolaterally adjacent to the pedicle and impinge on the descending root. In cervical regions of the vertebral column, cervical disc protrusions often become ossified and are termed disc osteophyte bars. Figure 2.34 disc protrusion. T2 weighted magnetic resonance images of the lumbar region of the vertebral column. A. Sagittal plane. B. Axial plane. In the clinic, joint diseases. Some diseases have a predilection for synovial joints rather than symphyses. A typical example is rheumatoid arthritis, which primarily affects synovial joints and synovial bursae, resulting in destruction of the joint and its lining. Symphyses are usually preserved. Ligaments. Joints between vertebrae are reinforced and supported by numerous ligaments, which pass between vertebral bodies and interconnect components of the vertebral arches. Anterior and posterior longitudinal ligaments. The anterior and posterior longitudinal ligaments are on the anterior and posterior surfaces of the vertebral bodies and extend along most of the vertebral column. Figure 2.35. The anterior longitudinal ligament is attached superiorly to the base of the skull and extends inferiorly to attach to the anterior surface of the sacrum. Along its length, it is attached to the vertebral bodies and intervertebral discs. The posterior longitudinal ligament is on the posterior surfaces of the vertebral bodies and lines the anterior surface of the vertebral canal. Like the anterior longitudinal ligament, it is attached along its length to the vertebral bodies and intervertebral discs. The upper part of the posterior longitudinal ligament that connects CII to the intracranial aspect of the base of the skull is termed the tectorial membrane. See figure 2.20b. Ligamenta flava. The ligamenta flava on each side pass between the laminae of adjacent vertebrae. Figure 2.36. These thin, broad ligaments consist predominantly of elastic tissue and form part of the posterior surface of the vertebra. Figure 2.35 anterior and posterior longitudinal ligaments of vertebral column canal. Each ligamentum flavum runs between the posterior surface of the lamina on the vertebra below to the anterior surface of the lamina of the vertebra above. The ligamenta flava resist separation of the laminae in flexion and assist in extension back to the anatomical position, supraspinous ligament and ligamentum nuchae. The supraspinous ligament connects and passes along the tips of the vertebral spinous processes from vertebra CVI to the sacrum. Figure 2.37. From vertebra CVII to the skull, the ligament becomes structurally distinct from more caudal parts of the ligament and is called the ligamentum nuchae. The ligamentum nuchae is a triangular sheet-like structure in the median sagittal plane. The base of the triangle is attached to the skull from the external occipital protuberance to the foramen magnum, and the apex is attached to the tip of the spinous process of vertebra CVII. The deep side of the triangle is attached to the posterior tubercle of vertebra CI and the spinous processes of the other cervical vertebrae. The ligamentum nuchii supports the head. It resists flexion and facilitates returning the head to the anatomical position. The broad lateral surfaces and the posterior edge of the ligament provide attachment for adjacent muscles, interspinous ligaments. Interspinous ligaments pass between adjacent vertebral spinous processes, figure 2.38. They attach from the base to the apex of each spinous process and blend with the supraspinous ligament posteriorly and the ligamenta flava anteriorly on each side. Figure 2.37 supraspinous ligament and ligamentum nuchii. Figure 2.38 interspinous ligaments. In the clinic, vertebral fractures. Vertebral fractures can occur anywhere along the vertebral column. In most instances, the fracture will heal under appropriate circumstances. At the time of injury, it is not the fracture itself, but related damage to the contents of the vertebral canal and the surrounding tissues that determines the severity of the patient's condition. Vertebral column stability is divided into three arbitrary clinical columns. The anterior column consists of the vertebral bodies and the anterior longitudinal ligament. The middle column comprises the vertebral body and the posterior longitudinal ligament, and the posterior column is made up of the ligamenta flava, interspinous ligaments, supraspinous ligaments, and the ligamentum nuchii in the cervical vertebral column. Destruction of one of the clinical columns is usually a stable injury requiring little more than rest and appropriate. In the clinic, ligamenta flava. The ligamenta flava are important structures associated with the vertebral canal. Figure 2.39. In degenerative conditions of the vertebral column, the ligamenta flava may hypertrophy. This is often associated with hypertrophy and arthritic change of the zygapophyseal joints. In combination, zygapophyseal joint hypertrophy, ligamenta flava hypertrophy, and a mild disc protrusion can reduce the dimensions of the vertebral canal, producing the syndrome of spinal stenosis. Figure 2.39 axial slice MRI through the lumbar spine demonstrating bilateral hypertrophy of the ligamentum flavum. Analgesia, disruption of two columns, is highly likely to be unstable and requires fixation and immobilization. A three-column spinal injury usually results in a significant neurological event and requires fixation to prevent further extension of the neurological defect and to create vertebral column stability. At the craniocervical junction, a complex series of ligaments create stability. If the traumatic incident disrupts craniocervical stability, the chances of a significant spinal cord injury are extremely high. The consequences are quadriplegia. In addition, respiratory function may be compromised by paralysis of the phrenic nerve, which arises from spinal nerves C3 to C5, and severe hypotension, low blood pressure may result from central disruption of the sympathetic part of the autonomic division of the nervous system. Continues. In the clinic, Kant, mid and lower cervical vertebral column disruption may produce a range of complex neurological problems involving the upper and lower limbs. Although below the level of C5, respiratory function is unlikely to be compromised. Lumbar vertebral column injuries are rare. When they occur, they usually involve significant force. Knowing that a significant force is required to fracture a vertebra, one must assess the abdominal organs and the rest of the axial skeleton for further fractures and visceral rupture. Vertebral injuries may also involve the soft tissues and supporting structures between the vertebrae. Typical examples of this are the unifacetal and bifacetal cervical vertebral dislocations that occur in hyperflexion injuries, pars interarticularis fractures. The pars interarticularis is a clinical term to describe the specific region of a vertebra between the superior and inferior facet zygapophyseal joints, figure 2.40a. This region is susceptible to trauma, especially in athletes. If a fracture occurs around the pars interarticularis, the vertebral body may slip anteriorly and compress the vertebral canal. The most common sites for pars interarticularis fractures are the LIV and LV levels. Figure 2.40 BC. Clinicians often refer to parts of the back in shorthand, terms that are not strictly anatomical. For example, facet. Joints and apophyseal joints are terms used instead of zygapophyseal joints, and spinal column is used instead of vertebral column. It is possible for a vertebra to slip anteriorly upon its inferior counterpart without a pars interarticularis fracture. Usually this is related to abnormal anatomy of the facet joints, facet joint degenerative change. This disorder is termed spondylolisthesis. Figure 2.40 radiograph of lumbar region of vertebral column, oblique view, Scotty dog. A normal radiograph of lumbar region of vertebral column, oblique view. In this view, the transverse process nose, pedicle eye, superior articular process ear, inferior articular process front leg, and pars interarticularis neck resemble a dog. A fracture of the pars interarticularis is visible as a break in the neck of the dog, or the appearance of a collar. B. Fracture of pars interarticularis. C. CT of lumbar spine shows fracture of the LV pars interarticularis. In the clinic, surgical procedures on the back, discectomy, laminectomy, a prolapsed intervertebral disc may impinge upon the meningeal thecal sac cord and most commonly the nerve root, producing symptoms attributable to that level. In some instances, the disc protrusion will undergo a degree of involution that may allow symptoms to resolve without intervention. In some instances, pain, loss of function, and failure to resolve may require surgery to remove the disc protrusion. It is of the utmost importance that the level of the disc protrusion is identified before surgery. This may require MRI scanning and on-table fluoroscopy to prevent operating on the wrong level. A midline approach to the right or to the left of the spinous processes will depend upon the most prominent site of the disc bulge. In some instances, removal of the lamina will increase the potential space and may relieve symptoms. Some surgeons perform a small fenestration windowing within the ligamentum flavum. This provides access to the canal. The meningeal sac and its contents are gently retracted, exposing the nerve root and the offending disc. The disc is dissected free, removing its effect on the nerve root and the canal. Spinal fusion. Spinal fusion is performed when it is necessary to fuse one vertebra with the corresponding superior or inferior vertebra, and in some instances, multi-level fusion may be necessary. Indications are varied, though they include stabilization after fracture, stabilization related to tumor infiltration, and stabilization when mechanical pain is produced either from the disc or from the posterior elements. There are a number of surgical methods in which a fusion can be performed through either a posterior approach infusing the posterior elements, an anterior approach by removal of the disc and either disc replacement or anterior fusion, or in some instances, a 360-degree fusion where the posterior elements and the vertebral bodies are fused. Figure 2.4 1AB. Figure 2.4 1A anterior lumbar interbody fusion Aleph. B. Posterior lumbar interbody fusion Plif. Back musculature. Muscles of the back are organized into superficial, intermediate, and deep groups. Muscles in the superficial and intermediate groups are extrinsic muscles because they originate embryologically from locations other than the back. They are innervated by anterior rami of spinal nerves when a superficial group consists of muscles related to and involved in movements of the upper limb. When 10, the intermediate group consists of muscles attached to the ribs and may serve a respiratory function. Muscles of the deep group are intrinsic muscles because they develop in the back. They are innervated by a posterior rami of spinal nerves and are directly related to movements of the vertebral column and head, superficial group of back muscles. The muscles in the superficial group are immediately deep to the skin and superficial fascia, figs, 2.42 to 2.45. They attach the superior part of the appendicular skeleton, clavicle, scapula, and humerus to the axial skeleton, skull, ribs, and vertebral column. Because these muscles are primarily involved with movements of this part of the appendicular skeleton, they are sometimes referred to as the appendicular group. Muscles in the superficial group include the trapezius, latissimus dorsi, rhomboid major, rhomboid minor, and levator scapulae. The rhomboid major, rhomboid minor, and levator scapulae muscles are located deep to the trapezius muscle in the superior part of the back. Figure 2.4. Two superficial group of back muscles, trapezius and latissimus dorsi. Figure 2.43. Superficial group of back muscles, trapezius and latissimus dorsi, with rhomboid major, rhomboid minor, and levator scapulae located deep to trapezius in the superior part of the back, trapezius. Each trapezius muscle is flat and triangular, with the base of the triangle situated along the vertebral column, the muscle's origin, and the apex pointing toward the tip of the shoulder. The muscle's insertion, figure 2.43 in table 2.1. The muscles on both sides together form a trapezoid. The superior fibers of the trapezius, from the skull and upper portion of the vertebral column, descend to attach to the lateral third of the clavicle and to the acromion of the scapula. Contraction of these fibers elevates the scapula. In addition, the superior and inferior fibers work together to rotate the lateral aspect of the scapula upward, which needs to occur when raising the upper limb above the head. Motor innervation of the trapezius is by the accessory nerve Xi, which descends from the neck onto the deep surface of the muscle, figure 2.44. Proprioceptive fibers from the trapezius pass in the branches of the cervical plexus and enter the spinal cord at spinal cord levels C3 and C4. The blood supply to the trapezius is from the superficial branch of the transverse cervical artery, the acromial branch of the suprascapular artery, and the dorsal branches of posterior intercostal arteries. Figure 2.4. 5 rhomboid muscles and levator scapulae, table 2.1. Superficial appendicular group of back muscles, muscle trapezius, latissimus dorsi, levator scapulae, rhomboid major, rhomboid minor origin, superior nuchal line, external occipital, protuberance, ligamentum nuchae, spinous processes of CVII to texii, spinous processes of TVII to LV and sacrum, iliac crest, ribs X to ixi, transverse processes of CI to civ, spinous processes of TI to TV, lower portion of ligamentum nuchae, spinous processes of CVII and TI insertion, lateral 1/3 of clavicle, acromion, spine of scapula floor, of intertubercular sulcus of humerus upper portion, medial border of scapula, medial border of scapula between spine and inferior angle, medial border of scapula at spine of scapula innervation motor, accessory nerve, Xi, proprioception, C3 and C4, thoracodorsal nerve, C6 to C8, C3 to C4, and dorsal scapular nerve, C4, C5, dorsal scapular nerve, C4, C5, dorsal scapular nerve, C4, C5 function assists in rotating the scapula during abduction of humerus above horizontal. Upper fibers elevate, middle fibers adduct, and lower fibers depress scapula extends, adducts, and medially rotates humerus, elevates scapula retracts adducts, and elevates scapula retracts adducts, and elevates scapula. Latissimus dorsi. Latissimus dorsi is a large, flat, triangular muscle that begins in the lower portion of the back and tapers as it ascends to a narrow tendon that attaches to the humerus anteriorly, figs 2.42 to 2.45, and table 2.1. As a result, movements associated with this muscle include extension, adduction, and medial rotation of the upper limb. The latissimus dorsi can also depress the shoulder, preventing its upward movement. The thoracodorsal nerve of the brachial plexus innervates the latissimus dorsi muscle. Associated with this nerve is the thoracodorsal artery, which is the primary blood supply of the muscle. Additional small arteries come from dorsal branches of posterior intercostal and lumbar arteries. Levator scapulae. Levator scapulae is a slender muscle that descends from the transverse processes of the upper cervical vertebrae to the upper portion of the scapula on its medial border at the superior angle figs 2.43 and 2.45 and table 2.1. It elevates the scapula and may assist other muscles in rotating the lateral aspect of the scapula inferiorly. The levator scapulae is innervated by branches from the anterior rami of spinal nerves C3 and C4, and the dorsal scapular nerve, and its arterial supply consists of branches primarily from the transverse and ascending cervical arteries, rhomboid minor and rhomboid major. The two rhomboid muscles are inferior to levator scapulae, figure 2.45 and table 2.1. Rhomboid minor is superior to rhomboid major, and is a small cylindrical muscle that arises from the ligamentum nuchae of the neck and the spinous processes of vertebrae CVI and TI, and attaches to the medial scapular border opposite the root of the spine of the scapula. The larger rhomboid major originates from the spinous processes of the upper thoracic vertebrae and attaches to the medial scapular border inferior to rhomboid minor. The two rhomboid muscles work together to retract or pull the scapula toward the vertebral column. With other muscles, they may also rotate the lateral aspect of the scapula inferiorly. The dorsal scapular nerve, a branch of the brachial plexus, innervates both rhomboid muscles, figure 2.46. Intermediate group of back muscles. The muscles in the intermediate group of back muscles consist of two thin muscular sheets in the superior and inferior regions of the back, immediately deep to the muscles in the superficial group, figure 2.47 and table 2.2. Fibers from these two serratus posterior muscles, serratus posterior superior and serratus posterior inferior, pass obliquely outward from the vertebral column to attach to the ribs. This positioning suggests a respiratory function, and at times these muscles have been referred to as the respiratory group. Serratus posterior superior is deep to the rhomboid muscles, whereas serratus posterior inferior is deep to the latissimus dorsi. Both serratus posterior muscles are attached to the vertebral column and associated structures medially, and either descend the fibers of the serratus posterior superior or ascend the fibers of the serratus posterior inferior to attach to the ribs. These two muscles therefore elevate and depress the ribs. The serratus posterior muscles are innervated by segmental branches of anterior rami of intercostal nerves. Their vascular supply is provided by a similar segmental pattern through the intercostal arteries. Figure 2.47, table 2.2, intermediate respiratory group of back muscles. Muscle serratus posterior superior, serratus posterior inferior origin. Lower portion of ligamentum nuchae, spinous processes of CVII to TII, and supraspinous ligaments, spinous processes of TXI to LI, and supraspinous ligaments insertion. Upper border of ribs 2 to V, just lateral to their angles, lower border of ribs 9 to Schwi, just lateral to their angles, innervation. Anterior rami of upper thoracic nerves, 2 to T5, anterior rami of lower thoracic nerves. 9 to T12 function elevates ribs 2 to V, depresses ribs 9 to squat, and may prevent lower ribs from being elevated when the diaphragm contracts. Deep group of back muscles. The deep or intrinsic muscles of the back extend from the pelvis to the skull and are innervated by segmental branches of the posterior rami of spinal nerves. They include the extensors and rotators of the head and neck, the splenius capitis and cervicis spinotransversalis muscles, the extensors and rotators of the vertebral column, the erector spinae and transversalis spinalis and band, the short segmental muscles, the interspinalis and intertransversari, The vascular supply to this deep group of muscles is through branches of the vertebral, deep cervical, occipital, transverse cervical, posterior intercostal, subcostal, lumbar, and lateral sacral arteries, thoracolumbar fascia. The thoracolumbar fascia covers the deep muscles of the back and trunk, figure 2.48. This fascial layer is critical to the overall organization and integrity of the region. Superiorly, it passes anteriorly to the serratus posterior muscle and is continuous with deep fascia in the neck. In the thoracic region, it covers the deep muscles and separates them from the muscles in the superficial and intermediate groups. Medially, it attaches to the spinous processes of the thoracic vertebrae and, laterally, to the angles of the ribs. The medial attachments of the latissimus dorsi and serratus posterior inferior muscles blend into the thoracolumbar fascia. In the lumbar region, the thoracolumbar fascia consists of 3 layers. The posterior layer is thick and is attached to the spinous processes of the lumbar vertebrae and sacral vertebrae and to the supraspinous ligament. From these attachments, it extends laterally to cover the erector spinae. The middle layer is attached medially to the tips of the transverse processes of the lumbar vertebrae and intertransverse ligaments. Inferiorly, it is attached to the iliac crest and superiorly to the lower border of rib 12. The anterior layer covers the anterior surface of the quadratus lumborum muscle, a muscle of the posterior abdominal wall, and is attached medially to the transverse processes of the lumbar vertebrae. Inferiorly, it is attached to the iliac crest, and superiorly, it forms the lateral arcuate ligament for attachment of the diaphragm. The posterior and middle layers of the thoracolumbar fascia come together at the lateral margin of the erector spinae, figure 2.48, at the lateral border of the quadratus lumborum. The anterior layer joins them and forms the aponeurotic origin for the transversus abdominis muscle of the abdominal wall. Spinotransversalis muscles. The 2 spinotransversalis muscles run from the spinous processes and ligamentum nuchae upward and laterally, figure 2.49 and table 2.3. The splenius capitis is a broad muscle attached to the occipital bone and mastoid process of the temporal bone. In the splenius cervicis is a narrow muscle attached to the transverse processes of the upper cervical vertebrae. Together, the spinotransversalis muscles draw the head backward, extending the neck. Individually, each muscle rotates the head to one side, the same side as the contracting muscle. Figure 2.4. 9 deep group of back muscles, spinotransversalis muscles, splenius capitis and splenius cervicis. Table 2.3, spinotransversalis muscles, muscle splenius, capitis, splenius, cervicis origin, lower half of ligamentum nuchae, spinous processes of CVII to TIV, spinous processes of TI to TVI, insertion mastoid process, skull below lateral 1/3 of superior, nuchal line transverse processes of CI to CII, innervation posterior rami of middle, cervical nerves posterior rami of lower cervical nerves function together. Draw head backward, extending neck individually. Draw and rotate head to one side. Turn face to same side together. Extend neck individually. Draw and rotate head to one side. Turn face to same side. Erector spinae muscles. The erector spinae is the largest group of intrinsic back muscles. The muscles lie posterolaterally to the vertebral column, between the spinous processes medially and the angles of the ribs laterally. They are covered in the thoracic and lumbar regions by thoracolumbar fascia and the serratus posterior, inferior rhomboid, and splenius muscles. The mass arises from a broad, thick tendon attached to the sacrum, the spinous processes of the lumbar and lower thoracic vertebrae, and the iliac crest, figure 2.50 and table 2.4. It divides in the upper lumbar region into 3 vertical columns of muscle, each of which is further subdivided regionally: lumborum, thoracis, cervicis, and capitis, depending on where the muscles attach superiorly. Figure 2.50, deep group of back muscles, erector spinae muscles. Table 2.4, erector spinae group of back muscles. Muscle origin insertion. Iliocostalis, lumborum sacrum. Spinous processes of lumbar and lower two angles of the lower 6 or 7 ribs thoracic vertebrae and their supraspinous ligaments, and the iliac crest iliocostalis thoracis angles of the lower 6 ribs angles of the upper 6 ribs, and the transverse process of CVII iliocostalis cervicis angles of ribs 2 to vi. Transverse processes of Siftus CVI longissimus thoracis blends with iliocostalis in lumbar region and is transverse processes of all thoracic vertebrae and just attached to transverse processes of lumbar vertebrae lateral to the tubercles of the lower 9 or 10 ribs. Longissimus cervicis, transverse processes of upper 4 or 5 thoracic, transverse processes of CII to CVI vertebrae longissimus capitis, transverse processes of upper 4 or 5 thoracic posterior margin of the mastoid process vertebrae, and articular processes of lower 3 or 4 cervical vertebrae spinalis thoracis spinous processes of TX or TXI to lie spinous processes of TI to TVII. Varies spinalis cervicis, lower part of ligamentum nuchae and spinous process. Spinous process of CII, axis of CVII, sometimes TI to TI. Spinalis capitis usually blends with semispinalis capitis with semispinalis capitis. The outer or most laterally placed column of the erector spinae muscles is the iliocostalis, which is associated with the costal elements and passes from the common tendon of origin to multiple insertions into the angles of the ribs and the transverse processes of the lower cervical vertebrae. The middle or intermediate column is the longissimus, which is the largest of the erector spinae subdivision extending from the common tendon of origin to the base of the skull. Throughout this vast expanse, the lateral positioning of the longissimus muscle is in the area of the transverse processes of the various vertebrae. The most medial muscle column is the spinalis, which is the smallest of the subdivisions and interconnects the spinous processes of adjacent vertebrae. The spinalis is most constant in the thoracic region and is generally absent in the cervical region. It is associated with a deeper muscle, the semispinalis capitis, as the erector spinae group approaches the skull. The muscles in the erector spinae group are the primary extensors of the vertebral column and head. Acting bilaterally, they straighten the back, returning it to the upright position from a flexed position, and pull the head posteriorly. They also participate in controlling vertebral column flexion by contracting and relaxing in a coordinated fashion. Acting unilaterally, they bend the vertebral column laterally. In addition, unilateral contractions of muscles attached to the head turn the head to the actively contracting side. Transversospinalis muscles. The transversospinalis muscles run obliquely upward and medially from transverse processes to spinous processes, filling the groove between these two vertebral projections, figure 2.51 and table 2.5. They are deep to the erector spinae and consist of 3 major subgroups: the semispinalis, multifidus, and rotatoris muscles. The semispinalis muscles are the most superficial collection of muscle fibers in the transversospinalis group. These muscles begin in the lower thoracic region and end by attaching to the skull, crossing between 4 and 6 vertebrae from their point of origin to point of attachment. Semispinalis muscles are found in the thoracic and cervical regions and attached to the occipital bone at the base of the skull. On deep to the semispinalis is the second group of muscles, the multifidus. Muscles in this group span the length of the vertebral column, passing from a lateral point of origin upward and medially to attach to spinous processes and spanning between 2 and 4 vertebrae. The multifidus muscles are present throughout the length of the vertebral column but are best developed in the lumbar region. The small rotatoris muscles are the deepest of the transversospinalis group. They are present throughout the length of the vertebral column but are best developed in the thoracic region. Their fibers pass upward immediately from transverse processes to spinous processes, crossing 2 vertebrae long rotators or attaching to an adjacent vertebra short rotators. Figure 2.5. One deep group of back muscles, transverse spinalis and segmental muscles. Table 2.5 transverse spinalis group of back muscles. Muscle origin, insertion, semispinalis, thoracis, transverse processes of TVI to TX, spinous processes of upper 4 thoracic and lower. 2 cervical vertebrae, semispinalis, cervicis, transverse processes of upper 5 or 6 thoracic vertebrae, spinous processes of CII axis. To CV, semispinalis capitis, transverse processes of TI to TVI or TVII and CVII and medial area. Between the superior and inferior articular processes of CV to CVI nuchal lines of occipital bone. Multifidus sacrum, origin of erector spinae, posterior superior iliac base of spinous processes of all vertebrae from spine. Mammillary processes of lumbar vertebrae, transverse LV to CII axis processes of thoracic vertebrae, and articular processes of lower 4 cervical vertebrae rotatores, lumborum transverse processes of lumbar vertebrae, spinous processes of lumbar vertebrae, rotatores, thoracis transverse processes of thoracic vertebrae, spinous processes of thoracic vertebrae, rotatores, cervices, articular processes of cervical vertebrae, spinous processes of cervical vertebrae. When muscles in the transversal spinalis group contract bilaterally, they extend the vertebral column, an action similar to that of the erector spinae group. However, when muscles on only one side contract, they pull the spinous processes toward the transverse processes on that side, causing the trunk to turn or rotate in the opposite direction. One muscle in the transversal spinalis group, the semispinalis capitis, has a unique action because it attaches to the skull. Contracting bilaterally, this muscle pulls the head posteriorly, whereas unilateral contraction pulls the head posteriorly and turns it, causing the chin to move superiorly and turn toward the side of the contracting muscle. These actions are similar to those of the upper erector spinae, segmental muscles. The 2 groups of segmental muscles, figure 2.51 and table 2.6, are deeply placed in the back and innervated by posterior rami of spinal nerves. The first group of segmental muscles are the levator costorum muscles, which arise from the transverse processes of vertebrae CVII and TI to TXI. They have an oblique, lateral, and downward direction and insert into the rib below the vertebra of origin in the area of the tubercle. Contraction elevates the ribs. The second group of segmental muscles are the true segmental muscles of the back, the interspinales, which pass between adjacent spinous processes, and the intertransversari, which pass between adjacent transverse processes. These postural muscles stabilize adjoining vertebrae during movements of the vertebral column to allow more effective action of the large muscle groups. Suboccipital muscles, a small group of deep muscles in the upper cervical region at the base of the occipital bone, move the head. They connect vertebra CI, the atlas, to vertebra C, the axis, and connect both vertebrae to the base of the skull. Because of their location, they are sometimes referred to as suboccipital muscles, FIGs. Be include in table 2.7. They include on each side muscle levatores costorum interspinalis intertransversari origin, short paired muscles arising from transverse processes of CVII to TXI, short paired muscles attached to the spinous processes of contiguous vertebrae, one on each side of the interspinous ligament, small muscles between the transverse processes of contiguous vertebrae insertion. The rib below vertebra of origin near tubercle function contraction elevates rib postural muscles that stabilize adjoining vertebrae during movements of vertebral column, postural muscles that stabilize adjoining vertebrae during movements of vertebral column. Figure 2.5. 2 deep group of back muscles, suboccipital muscles. This also shows the borders of the suboccipital triangle. Table 2.7 suboccipital group of back muscles, muscle rectus capitis posterior. major rectus capitis posterior, minor obliquus capitis superior, obliquus capitis inferior, origin spinous process of axis CII posterior, tubercle of atlas CI transverse process, of atlas CI spinous process of axis CII insertion, lateral portion occipital bone below inferior nuchal line, medial portion of occipital bone below inferior nuchal line occipital bone, between superior and inferior nuchal lines, transverse process of atlas CI, innervation posterior ramus of C1, posterior ramus of C1, posterior ramus of C1, posterior ramus of C1, function extension of head, rotation of face to same side as muscle extension of head, and bends it to same side rotation of face to same side. Rectus capitis posterior major, and rectus capitis posterior minor. Obliquus capitis inferior and obliquus capitis superior. Contraction of the suboccipital muscles extends and rotates the head at the atlanto-occipital and atlantoaxial joints respectively. The suboccipital muscles are innervated by the posterior ramus of the first cervical nerve, which enters the area between the vertebral artery and the posterior arch of the atlas, figure 2.52. The vascular supply to the muscles in this area is from branches of the vertebral and occipital arteries. The suboccipital muscles form the boundaries of the suboccipital triangle, an area that contains several important structures, figure 2.52. The rectus capitis posterior major muscle forms the medial border of the triangle, and the obliquus capitis superior muscle forms the lateral border. The obliquus capitis inferior muscle forms the inferior border. The contents of the suboccipital triangle include posterior ramus of CI, vertebral artery, and veins. In the clinic, nerve injuries affecting superficial back muscles, weakness in the trapezius caused by an interruption of the accessory nerve G may appear as drooping of the shoulder, inability to raise the arm above the head because of impaired rotation of the scapula, or weakness in attempting to raise the shoulder, i.e., shrug the shoulder against resistance. A weakness in, or an inability to use, the latissimus dorsi resulting from an injury to the thoracodorsal nerve diminishes the capacity to pull the body upward while climbing or doing a pull-up. An injury to the dorsal scapular nerve, which innervates the rhomboids, may result in a lateral shift in the position of the scapula on the affected side, i.e., the normal position of the scapula is lost because of the affected muscle's inability to prevent antagonistic muscles from pulling the scapula laterally. Spinal cord. The spinal cord extends from the foramen magnum to approximately the level of the disc between vertebrae Lee and Lei in adults, although it can end as high as vertebra TXI or as low as the disc between vertebrae Lee and Lee, figure 2.53. In neonates, the spinal cord extends approximately to vertebra Lie, but can reach as low as vertebra Liv. The distal end of the cord, the conus medullaris, is cone-shaped, a fine filament of connective tissue. The pile part of the filum terminale continues inferiorly from the apex of the conus medullaris. The spinal cord is not uniform in diameter along its length. It has two major swellings or enlargements in regions associated with the origin of spinal nerves that innervate the upper and lower limbs. A cervical enlargement occurs in the region associated with the origins of spinal nerves C5 to T1, which innervate the upper limbs. A lumbosacral enlargement occurs in the region associated with the origins of spinal nerves L1 to S3, which innervate the lower limbs. The external surface of the spinal cord is marked by a number of fissures in Salshi figure 2.54. The anterior median fissure extends the length of the anterior surface. The posterior median sulcus extends along the posterior surface, and posterolateral sulcus on each side of the posterior surface marks where the posterior rootlets of spinal nerves enter the cord. Internally, the cord has a small central canal surrounded by gray and white matter. The gray matter is rich in nerve cell bodies, which form longitudinal columns along the cord, and in cross-section, these columns form a characteristic H-shaped appearance in the central regions of the cord. The white matter surrounds the gray matter and is rich in nerve cell processes, which form large bundles or tracts that ascend and descend in the cord to other spinal cord levels or carry information to and from the brain. Vasculature, arteries. The arterial supply to the spinal cord comes from two sources. Figure 2.55. It consists of Figure 2.55 spinal cord. Not all segmental spinal arteries are shown. Figure 2.55. Cont B. Segmental supply of spinal cord. Now longitudinally oriented vessels arising superior to the cervical portion of the cord, which descend on the surface of the cord, and feeder arteries that enter the vertebral canal through the intervertebral foramina. At every level, these feeder vessels, or segmental spinal arteries, arise predominantly from the vertebral and deep cervical arteries in the neck, the posterior intercostal arteries in the thorax, and the lumbar arteries in the abdomen. After entering an intervertebral foramen, the segmental spinal arteries give rise to anterior and posterior radicular arteries. Figure 2.55. This occurs at every vertebral level. The radicular arteries follow and supply the anterior and posterior roots. At various vertebral levels, the segmental spinal arteries also give off segmental medullary arteries. Figure 2.55. These vessels pass directly to the longitudinally oriented vessels, reinforcing these. The longitudinal vessels consist of a single anterior spinal artery, which originates within the cranial cavity as the union of two vessels that arise from the vertebral arteries. The resulting single anterior spinal artery passes inferiorly, approximately parallel to the anterior median fissure, along the surface of the spinal cord, and two posterior spinal arteries, which also originate in the cranial cavity, usually arising directly from a terminal branch of each vertebral artery, the posterior inferior cerebellar artery. The right and left posterior spinal arteries descend along the spinal cord, each as two branches that bracket the posterolateral sulcus and the connection of posterior roots with the spinal cord. The anterior and posterior spinal arteries are reinforced along their length by 8 to 10 segmental medullary arteries. Figure 2.55. The largest of these is the arteria radicularis magna, or the artery of Adamkiewicz. Figure 2.55. This vessel arises in the lower thoracic or upper lumbar region, usually on the left side, and reinforces the arterial supply to the lower portion of the spinal cord, including the lumbar enlargement. Veins that drain the spinal cord form a number of longitudinal channels. Figure 2.56. Two pairs of veins on each side bracket the connections of the posterior and anterior roots to the cord. One midline channel parallels the anterior median fissure. One midline channel passes along the posterior median sulcus. These longitudinal channels drain into an extensive internal vertebral plexus in the extradural epidural space of the vertebral canal, which then drains into segmentally arranged vessels that connect with major systemic veins, such as the azygos system in the thorax. The internal vertebral plexus also communicates with intracranial veins. In the clinic, decitis. The intervertebral discs are poorly vascularized, however. Infection within the bloodstream can spread to the discs from the terminal branches of the spinal arteries within the vertebral body end plates, which lie immediately adjacent to the discs. Figure 2.57. Common sources of infection include the lungs and urinary tract. Figure 2.57 MRI of the spine. There is decitus of the T10-T11 intervertebral disc with destruction of the adjacent end plates. There is also a prevertebral abscess and an epidural abscess which impinges the cord. In the clinic, paraplegia and tetraplegia. An injury to the spinal cord in the cervical portion of the vertebral column can lead to varying degrees of impairment of sensory and motor function. Paralysis in all four limbs, termed quadriplegia or tetraplegia. An injury in upper levels. In the clinic, Fractures of the atlas and axis. Fractures of vertebra CI, the atlas, and vertebra CI, the axis, can potentially lead to the worst types of spinal cord injury, including death and paralysis due to injury of the brainstem, which contains the cardiac and respiratory centers. The atlas is a closed ring with no vertebral body. Axial loading injuries, such as hitting the head while diving into shallow water, or hitting the head on the roof of a car in a motor vehicle accident, can cause a burst type of fracture where the ring breaks at more than one site, figure 2.58. The British neurosurgeon Geoffrey Jefferson first described this fracture pattern in 1920. So these types of fractures are often called Jefferson fractures. Fractures of the axis usually occur due to severe hyperextension and flexion, which can result in fracture of the tip of the dens, base of the dens, or through the body of the atlas. In judicial hangings, there is hyperextension and distraction injury causing fracture through the atlas pedicles and spondylolisthesis of C2 on C3. This type of fracture is often called a hangman's fracture. In many cases of upper neck injuries, even in the absence of fractures to the atlas or axis, there may be injury to the atlantoaxial ligaments, which can render the neck unstable and pose severe risk to the brainstem and upper spinal cord. Figure 2.58 CT at the level of CI demonstrates two breaks in the closed ring of the atlas following an axial loading injury of the cervical vertebral column can result in death because of loss of innervation to the diaphragm. An injury to the spinal cord below the level of TI can lead to varying degrees of impairment in motor and sensory function, paralysis in the lower limbs termed paraplegia. Meninges. Spinal dura mater. The spinal dura mater is the outermost meningeal membrane and is separated from the bones forming the vertebral canal by an extradural space, figure 2.59. Superiorly, it is continuous with the intermeningeal layer of cranial dura mater at the foramen magnum of the skull. Inferiorly, the dural sac dramatically narrows at the level of the lower border of vertebrae and forms an investing sheath for the pile part of the filum terminale of the spinal cord. This terminal cord-like extension of dura mater, the dural part of the filum terminale, attaches to the posterior surface of the vertebral bodies of the coccyx. As spinal nerves and their roots pass laterally, they are surrounded by tubular sleeves of dura mater, which merge with and become part of the outer covering epineurium of the nerves, arachnoid mater. The arachnoid mater is a thin, delicate membrane against, but not adherent to, the deep surface of the dura. Figure 2.5. It is separated from the pia mater by the subarachnoid space. The arachnoid mater ends at the level of vertebra C, see figure 2.53, subarachnoid space. The subarachnoid space between the arachnoid and pia mater contains CSF figure 2.59. The subarachnoid space around the spinal cord is continuous at the foramen magnum with the subarachnoid space surrounding the brain. Inferiorly, the subarachnoid space terminates at approximately the level of the lower border of vertebra CC figure 2.53. Delicate strands of tissue arachnoid trabeculi continuous with the arachnoid mater on one side and the pia mater on the other. They span the subarachnoid space and interconnect the two adjacent membranes. Large blood vessels are suspended in the subarachnoid space by similar strands of material, which expand over the vessels to form a continuous external coat. The subarachnoid space extends farther inferiorly than the spinal cord. The spinal cord ends at approximately the disc between vertebrae and lii, whereas the subarachnoid space extends to approximately the lower border of vertebra C, see figure 2.53. The subarachnoid space is largest in the region inferior to the terminal end of the spinal cord, where it surrounds the cauda equina. As a consequence, CSF can be withdrawn from the subarachnoid space in the lower lumbar region without endangering the spinal cord. Pia mater. The spinal pia mater is a vascular membrane that firmly adheres to the surface of the spinal cord, figure 2.59. It extends into the anterior median fissure and reflects as sleeve-like coatings onto posterior and anterior rootlets and roots as they cross the subarachnoid space. As the roots exit the space, the sleeve-like coatings reflect onto the arachnoid mater. On each side of the spinal cord, a longitudinally oriented sheet of pia mater, the denticulate ligament extends laterally from the cord toward the arachnoid and dura mater, figure 2.59. Medially, each denticulate ligament is attached to the spinal cord in a plane that lies between the origins of the posterior and anterior rootlets, and laterally, each denticulate ligament forms a series of triangular extensions along its free border, with the apex of each extension being anchored through the arachnoid meter to the dura mater. The lateral attachments of the denticulate ligaments generally occur between the exit points of adjacent posterior and anterior rootlets. The ligaments function to position the spinal cord in the center of the subarachnoid space. Arrangement of structures in the vertebral canal. The vertebral canal is bordered anteriorly by the bodies of the vertebrae, intervertebral discs, and posterior longitudinal ligament, figure 2.60, laterally on each side by the pedicles and intervertebral foramina, and os and posteriorly by the laminae and ligamentum flava, and in the median plane, the roots of the interspinous ligaments and vertebral spinous processes. Between the walls of the vertebral canal and the dural sac is an extradural space containing a vertebral plexus of veins embedded in fatty connective tissue. The vertebral spinous processes can be palpated through the skin in the midline, in thoracic and lumbar regions of the back. Between the skin and spinous processes is a layer of superficial fascia. In lumbar regions, the adjacent spinous processes and the associated laminae on either side of the midline do not overlap, resulting in gaps between adjacent vertebral arches. When carrying out a lumbar puncture spinal tap, the needle passes between adjacent vertebral spinous processes through the supraspinous and interspinous ligaments and enters the extradural space. The needle continues through the dura and arachnoid mater and enters the subarachnoid space, which contains CSF. In the clinic, lumbar cerebrospinal fluid tap, a lumbar tap puncture is carried out to obtain a sample of CSF for examination. In addition, passage of a needle or conduit into the subarachnoid space, CSF space, is used to inject antibiotics, chemotherapeutic agents, and anesthetics. The lumbar region is an ideal site to access the subarachnoid space because the spinal cord terminates around the level of the disc between vertebrae Lee and Lee in the adult. The subarachnoid space extends to the region of the lower border of the C vertebra. There is therefore a large CSF-filled space containing lumbar and sacral nerve roots, but no spinal cord. Depending on the clinician's preference, the patient is placed in the lateral or prone position. A needle is passed in the midline in between the spinous processes into the extradural space. Further advancement punctures the dura and arachnoid mater to enter the subarachnoid space. Most needles push the roots away from the tip without causing the patient any symptoms. Once the needle is in the subarachnoid space, fluid can be aspirated. In some situations, it is important to measure CSF pressure. Local anesthetics can be injected into the extradural space or the subarachnoid space to anesthetize the sacral and lumbar nerve roots. Such anesthesia is useful for operations on the pelvis and the legs, which can then be carried out without the need for general anesthesia. When procedures are carried out, the patient must be in the erect position and not lying on his or her side or in the head-down position. If a patient lies on his or her side, the anesthesia is likely to be unilateral. If the patient is placed in the head-down position, the anesthetic can pass cranially and potentially depress respiration. In some instances, anesthesiologists choose to carry out extradural anesthesia. A needle is placed through the skin, supraspinous ligament, interspinous ligament, and ligamentum flava into the areolar tissue and fat around the dura mater. Anesthetic agent is introduced and diffuses around the vertebral canal to anesthetize the exiting nerve roots and diffuse into the subarachnoid space. Spinal nerves. Each spinal nerve is connected to the spinal cord by posterior and anterior roots Figure 2.61. The posterior root contains the processes of sensory neurons carrying information to the CNS, the cell bodies of the sensory neurons, which are derived embryologically from neural crest cells, are clustered in a spinal ganglion at the distal end of the posterior root, usually in the intervertebral foramen. The anterior root contains motor nerve fibers, which carry signals away from the CNS. The cell bodies of the primary motor neurons are in anterior regions of the spinal cord. Immediately, the posterior and anterior roots divide into rootlets, which attach to the spinal cord. A spinal segment is the area of the spinal cord that gives rise to the posterior and anterior rootlets, which will form a single pair of spinal nerves. Laterally, the posterior and anterior roots on each side join to form a spinal nerve. Each spinal nerve divides, as it emerges from an intervertebral foramen, into two major branches, a small posterior ramus and a much larger anterior ramus, figure 2.61. The posterior rami innervate only intrinsic back muscles, the epaxial muscles, and an associated narrow strip of skin on the back. The anterior rami innervate most other skeletal muscles, the hypaxial muscles of the body, including those of the limbs and trunk, and most remaining areas of the skin, except for certain regions of the head. Fig. Near the point of division into anterior and posterior rami, each spinal nerve gives rise to 2 to 4 small recurrent meningeal cinevertebral nerves, see figure 2.59. These nerves re-enter the intervertebral foramen to supply dura, ligaments, intervertebral discs, and blood vessels. All major somatic plexuses, cervical, brachial, lumbar, and sacral, are formed by anterior rami. Because the spinal cord is much shorter than the vertebral column, the roots of spinal nerves become longer and pass more obliquely from the cervical to coccygeal regions of the vertebral canal, figure 2.62. In adults, the spinal cord terminates at a level approximately between vertebrae li and lii, but this can range between vertebra txii and the disc between vertebrae li and lii. Consequently, posterior and anterior roots, forming spinal nerves, emerging between vertebrae in the lower regions of the vertebral column, are connected to the spinal cord at higher vertebral levels. Below the end of the spinal cord, the posterior and anterior roots of lumbar, sacral, and coccygeal nerves pass inferiorly to reach their exit points from the vertebral canal. This terminal cluster of roots is the cauda equina. Nomenclature of spinal nerves. There are approximately 31 pairs of spinal nerves, figure 2.62, named according to their position with respect to associated vertebrae. 8 cervical nerves, C1 to C8, and 12 thoracic nerves, T1 to T12, and 5 lumbar nerves, L1 to L5, and 5 sacral nerves, S1 to S5. Coccygeal nerve company, the first cervical nerve, C1, emerges from the vertebral canal between the skull and vertebra CI, figure 2.63. Therefore, cervical nerves C2 to C7 also emerge from the vertebral canal above their respective vertebrae. Because there are only 7 cervical vertebrae, C8 emerges between vertebrae CVII and TI. As a consequence, all remaining spinal nerves beginning with T1 emerge from the vertebral canal below their respective vertebrae. In the clinic, herpes zoster. Herpes zoster is the virus that produces chickenpox in children. In some patients, the virus remains dormant in the cells of the spinal ganglia. Under certain circumstances, the virus becomes activated and travels along the neuronal bundles to the areas supplied by that nerve, the dermatome. A rash ensues, which is characteristically exquisitely painful. Importantly, this typical dermatomal distribution is characteristic of this disorder. Fig. 2.63 nomenclature of the spinal nerves. In the clinic, back pain, alternative explanations. Back pain is an extremely common condition affecting almost all individuals at some stage during their life. It is of key clinical importance to identify whether the back pain relates to the vertebral column and its attachments or relates to other structures. The failure to consider other potential structures that may produce back pain can lead to significant mortality and morbidity. Pain may refer to the back from a number of organs situated in the retroperitoneum. Pancreatic pain in particular refers to the back and may be associated with pancreatic cancer and pancreatitis. Renal pain, which may be produced by stones in the renal collecting system or renal tumors, also typically refers to the back. More often than not, this is usually unilateral. However, it can produce central. Posterior back pain, enlarged lymph nodes in the pre- and para-aortic region, may produce central posterior back pain and may be a sign of solid tumor malignancy, infection, or Hodgkin's lymphoma. An enlarging abdominal aortic aneurysm, may cause back pain as it enlarges without rupture. Therefore, it is critical to think of this structure as a potential cause of back pain because treatment will be life-saving. Moreover, a ruptured abdominal aortic aneurysm may also cause acute back pain in the first instance. In all patients, back pain requires careful assessment not only of the vertebral column but also of the chest and abdomen in order not to miss other important anatomical structures that may produce signs and symptoms radiating to the back. Surface anatomy, back surface anatomy. Surface features of the back are used to locate muscle groups for testing peripheral nerves, to determine regions of the vertebral column, and to estimate the approximate position of the inferior end of the spinal cord. They are also used to locate organs that occur posteriorly in the thorax and abdomen. Absence of lateral curvatures. When viewed from behind, the normal vertebral column has no lateral curvatures. The vertical skin furrow between muscle masses on either side of the midline is straight. Figure 2.64. Figure 2.64, normal appearance of the back. A in women, B in men, primary and secondary curvatures in the sagittal plane. When viewed from the side, the normal vertebral column has primary curvatures in the thoracic and sacral coccygeal regions and secondary curvatures in the cervical and lumbar regions. The primary curvatures are concave anteriorly. The secondary curvatures are concave posteriorly. Useful nonvertebral skeletal landmarks. A number of readily palpable bony features provide useful landmarks for defining muscles and for locating structures associated with the vertebral column. Among these features are the external occipital protuberance, the scapula, and the iliac crest, figure 2.66. The external occipital protuberance is palpable in the midline at the back of the head just superior to the hairline. The spine, medial border, and inferior angle of the scapula are often visible and are easily palpable. The iliac crest is palpable along its entire length. From the anterior superior iliac spine at the lower lateral margin of the anterior abdominal wall to the posterior superior iliac spine near the base of the back. The position of the posterior superior iliac spine is often visible as a sacral dimple just lateral to the midline. Figure 2.6. 5 normal curvatures of the vertebral column. Fig. 2.6. 6 back of a woman with major palpable bony landmarks indicated. How to identify specific vertebral spinous processes. Identification of vertebral spinous processes. Figure 2.67a can be used to differentiate between regions of the vertebral column and facilitate visualizing the position of deeper structures, such as the inferior ends of the spinal cord and subarachnoid space. The spinous process of vertebra CII can be identified through deep palpation as the most superior bony protuberance in the midline inferior to the skull. Most of the other spinous processes, except for that of vertebra CVI, are not readily palpable because they are obscured by soft tissue. Figure 2.6 the back with the positions of vertebral spinous processes and associated structures indicated. A in a man, B in a woman with neck flexed. The prominent CVI and TI vertebral spinous processes are labeled. C in a woman with neck flexed to accentuate the ligamentum nuchae. The spinous process of CVII is usually visible as a prominent eminence in the midline at the base of the neck Figure 2.67b, particularly when the neck is flexed. Extending between CVII and the external occipital protuberance of the skull is the ligamentum nuchae, which is readily apparent as a longitudinal ridge when the neck is flexed, figure 2.67c. Inferior to the spinous process of CVII is the spinous process of TI, which is also usually visible as a midline protuberance. Often it is more prominent than the spinous process of CVII, figure 2.67ab. The root of the spine of the scapula is at the same level as the spinous process of vertebra T, and the inferior angle of the scapula is level with the spinous process of vertebra TV, figure 2.67a. The spinous process of vertebra TXII is level with the midpoint of a vertical line between the inferior angle of the scapula and the iliac crest, figure 2.67a. A horizontal line between the highest point of the iliac crest on each side crosses through the spinous process of vertebra liv. The ili and LV vertebral spinous processes can be palpated above and below the liv spinous process, respectively, figure 2.67a. The sacral dimples that mark the position of the posterior superior iliac spine are level with the SI vertebral spinous process, figure 2.67a. The tip of the coccyx is palpable at the base of the vertebral column between the gluteal masses, figure 2.67a. The tips of the vertebral spinous processes do not always lie in the same horizontal plane as their corresponding vertebral bodies. In thoracic regions, the spinous processes are long and sharply sloped downward, so that their tips lie at the level of the vertebral body below. In other words, the tip of the TI vertebral spinous process lies at vertebral level T of. In lumbar and sacral regions, the spinous processes are generally shorter and less sloped than in thoracic regions, and their palpable tips more closely reflect the position of their corresponding vertebral bodies. As a consequence, the palpable end of the spinous process of vertebra liv lies at approximately the liv vertebral level. Visualizing the inferior ends of the spinal cord and subarachnoid space, the spinal cord does not occupy the entire length of the vertebral canal. Normally in adults, it terminates at the level of the disc between vertebrae li and lii. However, it may end as high as TXII or as low as the disc between vertebrae li and lii. The subarachnoid space ends at approximately the level of vertebra C, figure 2.68a. Figure 2.68 back with the ends of the spinal cord and subarachnoid space indicated. A. In a man, 118. Figure 2.68. Conta back with the ends of the spinal cord and subarachnoid space indicated. B. In a woman lying on her side in a fetal position, which accentuates the lumbar vertebral spinous processes and opens the spaces between adjacent vertebral arches. Cerebrospinal fluid can be withdrawn from the subarachnoid space in lower lumbar regions without endangering the spinal cord. Because the subarachnoid space can be accessed in the lower lumbar region without endangering the spinal cord, it is important to be able to identify the position of the lumbar vertebral spinous processes. The liv vertebral spinous process is level with a horizontal line between the highest points on the iliac crests. In the lumbar region, the palpable ends of the vertebral spinous processes lie opposite their corresponding vertebral bodies. The subarachnoid space can be accessed between vertebral levels lii and liv, and between liv and LV, without endangering the spinal cord, figure 2.68b. The subarachnoid space ends at vertebral level psi, which is level with the sacral dimples marking the posterior superior iliac spines, identifying major muscles. A number of intrinsic and extrinsic muscles of the back can readily be observed and palpated. The largest of these are the trapezius and latissimus dorsi muscles, figure 2.69a and 2.69 billions. Retracting the scapula toward the midline can accentuate the rhomboid muscles, figure 2.69c, which lie deep to the trapezius muscle. The erector spinae muscles are visible as two longitudinal columns separated by a furrow in the midline. Figure 2.69a, fig 2.69 back muscles, A, in a man with latissimus dorsi, trapezius, and erector spinae muscles outlined. Continued. Figure 2.69 back muscles. B, in a man with arms abducted to accentuate the lateral margins of the latissimus dorsi muscles. C, in a woman with scapulae externally rotated and forcibly retracted to accentuate the rhomboid muscles. Clinical cases. Case 1, cauda equina syndrome. A 50-year-old man was brought to the emergency department with severe lower back pain that had started several days ago. In the past 24 hours, he has had 2 episodes of fecal incontinence and inability to pass urine, and now reports numbness and weakness in both his legs. The attending physician performed a physical examination and found that the man had reduced strength during knee extension, and when dorsiflexing his feet and toes, he also had reduced reflexes in his knees and ankles, numbness in the perineal saddle region, as well as reduced anal sphincter tone. The patient's symptoms and physical examination findings raised serious concern for compression of multiple lumbar and sacral nerve roots in the spine, affecting both motor and sensory pathways. His reduced power in extending his knees and reduced knee reflexes was suggestive of compression of the L4 nerve roots. His reduced ability to dorsiflex his feet and toes was suggestive of compression of the L5 nerve roots. His reduced ankle reflexes was suggestive of compression of the S1 and S2 nerve roots, and his perineal numbness was suggestive of compression of the S3, S4, and S5 nerve roots. A diagnosis of cauda equina syndrome was made, and the patient was transferred for an urgent MRI scan, which confirmed the presence of a severely herniating L2 to 3 disc compressing the cauda equina, giving rise to the cauda equina syndrome, figure 2.70. The patient underwent surgical decompression of the cauda equina and made a full recovery. The collection of lumbar and sacral nerve roots beyond the conus medullaris has a horsetail-like appearance, from which it derives its name, cauda equina. Compression of the cauda equina may be caused by a herniating disc, as in this case, fracture fragments following traumatic injury, tumor, abscess, or severe degenerative stenosis of the central canal. Cauda equina syndrome is classed as a surgical emergency to prevent permanent and irreversible damage to the compressed nerve roots. Figure 2.70 MRI of the lumbar spine reveals posterior herniation of the L2 to 3 disc, resulting in compression of the cauda equina filaments. Case 2, cervical spinal cord injury. A 45-year-old man was involved in a serious car accident. On examination, he had a severe injury to the cervical region of his vertebral column with damage to the spinal cord. In fact, his breathing became erratic and stopped. If the cervical spinal cord injury is above the level of C5, breathing is likely to stop. The phrenic nerve takes origin from C3, C4, and C5 and supplies the diaphragm. Breathing may not cease immediately if the lesion is just below C5, but does so as the cord becomes edematous and damage progresses superiorly. In addition, some respiratory and ventilatory exchange may occur by using neck muscles plus the sternocleidomastoid and trapezius muscles, which are innervated by the accessory nerve Xi. The patient was unable to sense or move his upper and lower limbs. The patient has paralysis of the upper and lower limbs and is therefore quadriplegic. If breathing is unaffected, the lesion is below the level of C5 or at the level of C5. The nerve supply to the upper limbs is via the brachial plexus, which begins at the C5 level. The site of the spinal cord injury is at or above the C5 level. It is important to remember that although the cord has been transected in the cervical region, the cord below this level is intact. Reflex activity may therefore occur below the injury, but communication with the brain is lost. Case 3, psoas abscess. A 25-year-old woman complained of increasing lumbar back pain. Over the ensuing weeks, she was noted to have an enlarging lump in the right groin, which was mildly tender to touch. On direct questioning, the patient also complained of a productive cough with sputum containing mucus and blood, and she had a mild temperature. The chest radiograph revealed a cavitating apical lung mass, which explains the pulmonary history. Given the age of the patient, a primary lung cancer is unlikely. The hemoptysis, coughing up blood in the sputum, and the rest of the history suggests the patient has a lung infection. Given the chest radiographic findings of a cavity in the apex of the lung, a diagnosis of tuberculosis TB was made. This was confirmed by bronchoscopy and aspiration of pus, which was cultured. During the patient's pulmonary infection, the tuberculous bacillus had spread via the blood to vertebra lee. The bone destruction began in the cancellous bone of the vertebral body close to the intervertebral discs. This disease progressed and eroded into the intervertebral disc, which became infected. The disc was destroyed, and the infected disc material extruded around the disc anteriorly and passed into the psoas muscle sheath. This is not an uncommon finding for a tuberculous infection of the lumbar portion of the vertebral column. As the infection progressed, the pus spread within the psoas muscle sheath beneath the inguinal ligament to produce a hard mass in the groin. This is a typical finding for a psoas abscess. Fortunately for the patient, there was no evidence of any damage within the vertebral canal. The patient underwent a radiologically guided drainage of the psoas abscess and was treated for over 6 months with a long-term antibiotic regimen. She made an excellent recovery with no further symptoms, although the cavities within the lungs remained. It healed with sclerosis. Case 4, dissecting thoracic aneurysm. A 72-year-old fit and healthy man was brought to the emergency department with severe back pain beginning at the level of the shoulder blades and extending to the mid-lumbar region. The pain was of relatively acute onset and was continuous. The patient was able to walk to the gurney as he entered the ambulance. However, at the emergency department, the patient complained of inability to use both legs. The attending physician examined the back thoroughly and found no significant abnormality. He noted that there was reduced sensation in both legs, and there was virtually no power in extensor or flexor groups. The patient was tachycardic, which was believed to be due to pain, and the blood pressure obtained in the ambulance measured 120/80ths. It was noted that the patient's current blood pressure was 80/40 millimeters Hg. However, the patient did not complain of typical clinical symptoms of hypotension. On first inspection, it is difficult to add up these clinical symptoms and signs. In essence, we have a progressive paraplegia associated with severe back pain and an anomaly in blood pressure measurements which are not compatible with the clinical state of the patient. It was deduced that the blood pressure measurements were obtained in different arms and both were reassessed. The blood pressure measurements were true. In the right arm, the blood pressure measured 120/80ths mm Hg, and in the left arm, the blood pressure measured 80/40ths mm Hg. This would imply deficiency of blood to the left arm. The patient was transferred from the emergency department to the CT scanner, and a scan was performed that included the chest, abdomen, and pelvis. The CT scan demonstrated a dissecting thoracic aortic aneurysm. Aortic dissection occurs when the tunica intima and part of the tunica media of the wall of the aorta becomes separated from the remainder of the tunica media and the tunica adventitia of the aorta wall. This produces a false lumen. Blood passes not only in the true aortic lumen, but also through a small hole into the wall of the aorta and into the false lumen. It often re-enters the true aortic lumen. Continues, case 4, Kant, inferiorly. This produces 2 channels through which blood may flow. The process of the aortic dissection produces considerable pain for the patient and is usually of rapid onset. Typically, the pain is felt between the shoulder blades and radiating to the back, and although the pain is not from the back musculature or the vertebral column, careful consideration of structures other than the back should always be sought. The difference in the blood pressure between the 2 arms indicates the level at which the dissection has begun. The point of entry is proximal to the left subclavian artery. At this level, a small flap has been created, which limits the blood flow to the left upper limb, giving the low blood pressure recording. The brachiocephalic trunk has not been affected by the aortic dissection, and hence blood flow remains appropriate to the right upper limb. Case 5, sacral tumor. 55-year-old woman came to her physician with sensory alteration in the right gluteal buttock region and in the intergluteal natal cleft. Examination also demonstrated low-grade weakness of the muscles of the foot and subtle weakness of the extensor hallucis longus, extensor digitorum longus, and fibularis tertius on the right. The patient also complained of some mild pain symptoms posteriorly in the right gluteal region. A lesion was postulated in the left sacrum. Pain in the right sacroiliac region could easily be attributed to the sacroiliac joint, which is often very sensitive to pain, the weakness of the intrinsic muscles of the foot, and the extensor hallucis longus, extensor digitorum longus, and fibularis tertius muscles raises the possibility of an abnormality affecting the nerves exiting the sacrum and possibly the lumbosacral junction. The altered sensation around the gluteal region toward the anus would also support these anatomical localizing features. An X-ray was obtained of the pelvis. The X-ray appeared on first inspection unremarkable. However, the patient underwent further investigation, including CT and MRI, which demonstrated a large. The paraplegia was caused by ischemia to the spinal cord. The blood supply to the spinal cord is from a single anterior spinal artery and 2 posterior spinal arteries. These arteries are fed via segmental spinal arteries at every vertebral level. There are a number of reinforcing arteries, segmental medullary arteries along the length of the spinal cord, the largest of which is the artery of Adamkiewicz. This artery of Adamkiewicz, a segmental medullary artery, typically arises from the lower thoracic or upper lumbar region, and unfortunately during this patient's aortic dissection, the origin of this vessel was disrupted. This produces acute spinal cord ischemia and has produced the paraplegia in the patient. Unfortunately, the dissection extended, the aorta ruptured, and the patient succumbed. Destructive lesion involving the whole of the left sacrum, extending into the anterior sacral foramina at the S1, S2, and S3 levels. Interestingly, plain radiographs of the sacrum may often appear normal on first inspection, and further imaging should always be sought in patients with a suspected sacral abnormality. The lesion was expansile and lytic. Most bony metastases are typically non-expansile. They may well erode the bone, producing lytic type of lesions, or may become very sclerotic prostate metastases and breast metastases. From time to time, we see a mixed pattern of lytic and sclerotic. There are a number of uncommon instances in which certain metastases are expansile and lytic. These typically occur in renal metastases and may be seen in multiple myeloma. The anatomical importance of these specific tumors is that they often expand and impinge upon other structures. The expansile nature of this patient's tumor within the sacrum was the cause for compression of the sacral nerve roots, producing her symptoms. The patient underwent a course of radiotherapy, had the renal tumor excised, and is currently undergoing a course of chemoimmunotherapy. Conceptual overview, general description. The thorax is an irregularly shaped cylinder with a narrow opening superior thoracic aperture superiorly and a relatively large opening inferior thoracic aperture inferiorly, figure 3.1. The superior thoracic aperture is open, allowing continuity with the neck. The inferior thoracic aperture is closed by the diaphragm. The musculoskeletal wall of the thorax is flexible and consists of segmentally arranged vertebrae, ribs, and muscles, and the sternum. The thoracic cavity enclosed by the thoracic wall and the diaphragm is subdivided into 3 major compartments, a left and a right pleural cavity, each surrounding a lung, and the mediastinum, figure 3.1, thoracic wall and cavity. The mediastinum is a thick, flexible, soft tissue partition oriented longitudinally in a median sagittal position. It contains the heart, esophagus, trachea, major nerves, and major systemic blood vessels. The pleural cavities are completely separated from each other by the mediastinum. Therefore, abnormal events in one pleural cavity do not necessarily affect the other cavity. This also means that the mediastinum can be entered surgically without opening the pleural cavities. Another important feature of the pleural cavities is that they extend above the level of rib Y. The apex of each lung actually extends into the root of the neck. As a consequence, abnormal events in the root of the neck can involve the adjacent pleura and lung, and events in the adjacent pleura and lung can involve the root of the neck. Functions: breathing. One of the most important functions of the thorax is breathing. The thorax not only contains the lungs, but also provides the machinery necessary, the diaphragm, thoracic wall, and ribs, for effectively moving air into and out of the lungs. Up and down movements of the diaphragm and changes in the lateral and anterior dimensions of the thoracic wall caused by movements of the ribs alter the volume of the thoracic cavity and are key elements in breathing. Protection of vital organs. The thorax houses and protects the heart, lungs, and great vessels. Because of the upward dome shape of the diaphragm, the thoracic wall also offers protection to some important abdominal viscera. Much of the liver lies under the right dome of the diaphragm, and the stomach and spleen lie under the left. The posterior aspects of the superior poles of the kidneys lie on the diaphragm and are anterior to rib 12 on the right and to ribs G and Schwill on the left. Conduit. The mediastinum acts as a conduit for structures that pass completely through the thorax from one body region to another, and for structures that connect organs in the thorax to other body regions. The esophagus, vagus nerves, and thoracic duct pass through the mediastinum as they course between the abdomen and neck. The phrenic nerves, which originate in the neck, also pass through the mediastinum to penetrate and supply the diaphragm. Other structures such as the trachea, thoracic aorta, and superior vena cava course within the mediastinum en route to and from major visceral organs in the thorax. Component parts: thoracic wall. The thoracic wall consists of skeletal elements and muscles, figure 3.1. Posteriorly, it is made up of 12 thoracic vertebrae and their intervening intervertebral discs. Laterally, the wall is formed by ribs 12 on each side and 3 layers of flat muscles, which span the intercostal spaces between adjacent ribs, move the ribs, and provide support for the intercostal spaces. And anteriorly, the wall is made up of the sternum, which consists of the manubrium of sternum, body of sternum, and xiphoid process. The manubrium of sternum, angled posteriorly on the body of sternum at the manubriosternal joint, forms the sternal angle, which is a major surface landmark used by clinicians in performing physical examinations of the thorax. The anterior distal end of each rib is composed of costal cartilage, which contributes to the mobility and elasticity of the wall. All ribs articulate with thoracic vertebrae posteriorly. Most ribs, from rib 2 to 9, have 3 articulations with the vertebral column. The head of each rib articulates with the body of its own vertebra and with the body of the vertebra above figure 3.2. As these ribs curve posteriorly, each also articulates with the transverse process of its vertebra. Anteriorly, the costal cartilages of ribs 1 to 7 articulate with the sternum. The costal cartilages of ribs 7 to X articulate with the inferior margins of the costal cartilages above them. Ribs, Xi and Xia, are called floating ribs because they do not articulate with other ribs, costal cartilages, or the sternum. Their costal cartilages are small, only covering their tips. The skeletal framework of the thoracic wall provides extensive attachment sites for muscles of the neck, abdomen, back, and upper limbs. A number of these muscles attach to ribs and function as accessory respiratory muscles. Some of them also stabilize the position of the first and last ribs. Fig. 3.2. Superior thoracic aperture, completely surrounded by skeletal elements. The superior thoracic aperture consists of the body of vertebrae posteriorly, the medial margin of rib eye on each side, and the manubrium anteriorly. The superior margin of the manubrium is in approximately the same horizontal plane as the intervertebral disc between vertebrae T and TI. The first ribs slope inferiorly from their posterior articulation with vertebra TI to their anterior attachment to the manubrium. Consequently, the plane of the superior thoracic aperture is at an oblique angle, facing somewhat anteriorly. At the superior thoracic aperture, the superior aspects of the pleural cavities, which surround the lungs, lie on either side of the entrance to the mediastinum, figure 3.3. Structures that pass between the upper limb and thorax pass over rib Y and the superior part of the pleural cavity as they enter and leave the mediastinum. Structures that pass between the neck and head and the thorax pass more vertically through the superior thoracic aperture. Inferior thoracic aperture. The inferior thoracic aperture is large and expandable. Bone, cartilage, and ligaments form its margin, figure 3.4a. The inferior thoracic aperture is closed by the diaphragm, and structures passing between the abdomen and thorax pierce or pass posteriorly to the diaphragm. Skeletal elements of the inferior thoracic aperture are the body of vertebra texani posteriorly and ribs false, and the distal end of rib sheath posterolaterally, the distal cartilaginous ends of ribs 7 to X, which unite to form the costal margin anterolaterally, and when the xiphoid process anteriorly. The joint between the costal margin and sternum lies roughly in the same horizontal plane as the intervertebral disc between vertebrae Tix and TX. In other words, the posterior margin of the inferior thoracic aperture is inferior to the anterior margin. When viewed anteriorly, the inferior thoracic aperture is tilted superiorly. Diaphragm. The musculotendinous diaphragm seals the inferior thoracic aperture, figure 3.4b. Generally, muscle fibers of the diaphragm arise radially from the margins of the inferior thoracic aperture and converge into a large central tendon. Because of the oblique angle of the inferior thoracic aperture, the posterior attachment of the diaphragm is inferior to the anterior attachment. The diaphragm is not flat, rather. It balloons superiorly on both the right and left sides to form domes. The right dome is higher than the left, reaching as far as rib 5 as the diaphragm contracts. The height of the domes decreases and the volume of the thorax increases. The esophagus and inferior vena cava penetrate the diaphragm. The aorta passes posterior to the diaphragm. Mediastinum. The mediastinum is a thick midline partition that extends from the sternum anteriorly to the thoracic vertebrae posteriorly, and from the superior thoracic aperture to the inferior thoracic aperture. A horizontal plane passing through the sternal angle and the intervertebral disc between vertebrae TIV and TV separates the mediastinum into superior and inferior parts, figure 3.5. The inferior part is further subdivided by the pericardium, which encloses the pericardial cavity surrounding the heart. The pericardium and heart constitute the middle mediastinum. The anterior mediastinum lies between the sternum and the pericardium. The posterior mediastinum lies between the pericardium and thoracic vertebrae. Pleural cavities. The two pleural cavities are situated on either side of the mediastinum, figure 3.6. Each pleural cavity is completely lined by a mesothelial membrane called the pleura. During development, the lungs grow out of the mediastinum, becoming surrounded by the pleural cavities. As a result, the outer surface of each organ is covered by pleura. Each lung remains attached to the mediastinum by a root formed by the airway, pulmonary blood vessels, lymphatic tissues, and nerves. The pleura lining the walls of the cavity is the parietal pleura, whereas that reflected from the mediastinum at the roots and onto the surfaces of the lungs is the visceral pleura. Only a potential space normally exists between the visceral pleura covering lung and the parietal pleura lining the wall of the thoracic cavity. The lung does not completely fill the potential space of the pleural cavity, resulting in recesses which do not contain lung and are important for accommodating changes in lung volume during breathing. The costodiaphragmatic recess, which is the largest and clinically most important recess, lies inferiorly between the thoracic wall and diaphragm. Fig. 3.5 Subdivisions of the mediastinum. Figure 3.6 Relationship to other regions. Neck. The superior thoracic aperture opens directly into the root of the neck. Figure 3.7 The superior aspect of each pleural cavity extends approximately 2 to 3 centimeters above rib-y and the costal cartilage into the neck. Between these pleural extensions, major visceral structures pass between the neck and superior mediastinum. In the midline, the trachea lies immediately anterior to the esophagus. Major blood vessels and nerves pass in and out of the thorax at the superior thoracic aperture anteriorly and laterally to these structures. Upper limb, an axillary inlet, or gateway to the upper limb, lies on each side of the superior thoracic aperture. These two axillary inlets in the superior thoracic aperture communicate superiorly with the root of the neck, figure 3.7. Each axillary inlet is formed by the superior margin of the scapula posteriorly, the clavicle anteriorly, and the lateral margin of ribeye medially. The apex of each triangular inlet is directed laterally and is formed by the medial margin of the coracoid process, which extends anteriorly from the superior margin of the scapula. The base of the axillary inlet's triangular opening is the lateral margin of rib-eye. Large blood vessels passing between the axillary inlet and superior thoracic aperture do so by passing over rib-eye. Proximal parts of the brachial plexus also pass between the neck and upper limb by passing through the axillary inlet. Abdomen. The diaphragm separates the thorax from the abdomen. Structures that pass between the thorax and abdomen either penetrate the diaphragm or pass posteriorly to it. Figure 3.8. The inferior vena cava pierces the central tendon of the diaphragm to enter the right side of the mediastinum near vertebral level TVIA. The esophagus penetrates the muscular part of the diaphragm to leave the mediastinum and enter the abdomen just to the left of the midline at vertebral level TX. Fig. 3.8 Major structures passing between abdomen and thorax. Aorta passes posteriorly to the diaphragm at the midline at vertebral level TXI, and numerous other structures that pass between the thorax and abdomen pass through or posterior to the diaphragm. Breast. The breasts, consisting of mammary glands, superficial fascia, and overlying skin, are in the pectoral region on each side of the anterior thoracic wall. Figure 3.9. Vessels, lymphatics, and nerves associated with the breast are as follows, and branches from the internal thoracic arteries and veins perforate the anterior chest wall on each side of the sternum to supply anterior aspects of the thoracic wall. Those branches associated mainly with the second to fourth intercostal spaces also supply the anteromedial parts of each breast. Lymphatic vessels from the medial part of the breast accompany the perforating arteries and drain into the parasternal nodes on the deep surface of the thoracic wall, and vessels and lymphatics associated with lateral parts of the breast emerge from or drain into the axillary region of the upper limb. Lateral and anterior branches of the fourth to sixth intercostal nerves carry general sensation from the skin of the breast. Fig. 3.9 Right breast. Key features. Vertebral level TIV fifth. When working with patients, physicians use vertebral levels to determine the position of important anatomical structures within body regions. The horizontal plane passing through the disc that separates thoracic vertebrae TIV and TV is one of the most significant planes in the body, figure 3.10, because it passes through the sternal angle anteriorly, marking the position of the anterior articulation of the costal cartilage of rib 2 with the sternum. The sternal angle is used to find the position of rib 2 as a reference for counting ribs. Because of the overlying clavicle, ribeye is not palpable. Separates the superior mediastinum from the inferior mediastinum and marks the position of the superior limit of the pericardium. It marks where the arch of the aorta begins and ends, passes through the site where the superior vena cava penetrates the pericardium to enter the heart. One is the level at which the trachea bifurcates into right and left main bronchi and marks the superior limit of the pulmonary trunk. Venous shunts from left to right. The right atrium is a chamber of the heart that receives deoxygenated blood returning from the body. It lies on the right side of the midline, and the two major veins, the superior and inferior venae cavae, that drain into it are also located on the right side of the body. This means that to get to the right side of the body, all blood coming from the left side has to cross the midline. This left to right shunting is carried out by a number of important, and in some cases very large veins, several of which are in the thorax, figure 3.11. In adults, the left brachiocephalic vein crosses the midline immediately posterior to the manubrium and delivers blood from the left side of the head and neck, the left upper limb, and part of the left thoracic wall into the superior vena cava. The hemiazygos and accessory hemiazygos veins drain posterior and lateral parts of the left thoracic wall, pass immediately anterior to the bodies of thoracic vertebrae, and flow into the azygos vein on the right side, which ultimately connects with the superior vena cava. Segmental neurovascular supply of thoracic wall. The arrangement of vessels and nerves that supply the thoracic wall reflects the segmental organization of the wall. Arteries to the wall arise from two sources, a thoracic aorta, which is in the posterior mediastinum, and a pair of vessels, the internal thoracic arteries, which run along the deep aspect of the anterior thoracic wall on either side of the sternum. Posterior and anterior intercostal vessels branch segmentally from these arteries and pass laterally around the wall, mainly along the inferior margin of each rib, figure 3.12a. Running with these vessels are intercostal nerves, the anterior rami of thoracic spinal nerves, which innervate the wall, related parietal pleura, and associated, fig 3.12a. Segmental neurovascular supply of thoracic wall, figure 3.12. Cont B. Anterior view of thoracic dermatomes associated with thoracic spinal nerves. C. Lateral view of dermatomes associated with thoracic spinal nerves. Skin. The position of these nerves and vessels relative to the ribs must be considered when passing objects, such as chest tubes, through the thoracic wall. Dermatomes of the thorax generally reflect the segmental organization of the thoracic spinal nerves. Figure 3.12b. The exception occurs anteriorly and superiorly with the first thoracic dermatome, which is located mostly in the upper limb and not on the trunk. The anterior superior region of the trunk receives branches from the anterior ramus of C4 via supraclavicular branches of the cervical plexus. The highest thoracic dermatome on the anterior chest wall is T2, which also extends into the upper limb. In the midline, skin over the xiphoid process is innervated by T6. Dermatomes of T7 to T12 follow the contour of the ribs onto the anterior abdominal wall, figure 3.12c. Sympathetic system. All preganglionic nerve fibers of the sympathetic system are carried out of the spinal cord in spinal nerves, T1 to L2, figure 3.13. This means that sympathetic fibers found anywhere in the body ultimately emerge from the spinal cord as components of these spinal nerves. Preganglionic sympathetic fibers destined for the head are carried out of the spinal cord in spinal nerve T1, flexible wall, and inferior thoracic aperture. The thoracic wall is expandable because most ribs articulate with other components of the wall by true joints that allow movement, and because of the shape and orientation of the ribs, figure 3.14, a rib's posterior attachment is superior to its anterior attachment. Therefore, when a rib is elevated, it moves the anterior thoracic wall forward relative to the posterior wall, which is fixed. In addition, the middle part of each rib is inferior to its two ends, so that when this region of the rib is elevated, it expands the thoracic wall laterally. Finally, because the diaphragm is muscular, it changes the volume of the thorax in the vertical direction. Changes in the anterior, lateral, and vertical dimensions of the thoracic cavity are important for breathing. 138 figure 3.13 sympathetic trunks. Figure 3.1, 4 flexible thoracic wall and inferior thoracic aperture. Innervation of the diaphragm. The diaphragm is innervated by 2 phrenic nerves that originate, one on each side, as branches of the cervical plexus in the neck. Figure 3.15. They arise from the anterior rami of cervical nerves C3, C4, and C5, with the major contribution coming from C4. The phrenic nerves pass vertically through the neck, the superior thoracic aperture, and the mediastinum to supply motor innervation to the entire diaphragm, including the crura muscular extensions that attach the diaphragm to the upper lumbar vertebrae. In the mediastinum, the phrenic nerves pass anteriorly to the roots of the lungs. The tissues that initially give rise to the diaphragm are in an anterior position on the embryological disc before the head fold develops, which explains the cervical origin of the nerves that innervate the diaphragm. In other words, the tissue that gives rise to the diaphragm originates superior to the ultimate location of the diaphragm. Spinal cord injuries below the level of the origin of the phrenic nerve do not affect movement of the diaphragm. Fig. 3.15 Innervation of the diaphragm. Regional anatomy. The cylindrical thorax consists of, on a wall, 2 pleural cavities on one's end, the lungs and the mediastinum. The thorax houses the heart and lungs, acts as a conduit for structures passing between the neck and the abdomen, and plays a principal role in breathing. In addition, the thoracic wall protects the heart and lungs and provides support for the upper limbs. Muscles anchored to the anterior thoracic wall provide some of this support, and together with their associated connective tissues, nerves, and vessels, and the overlying skin and superficial fascia, define the pectoral region. Pectoral region. The pectoral region is external to the anterior thoracic wall and helps anchor the upper limb to the trunk. It consists of a superficial compartment containing skin, superficial fascia, and breasts, and a deep compartment containing muscles and associated structures. Nerves, vessels, and lymphatics in the superficial compartment emerge from the thoracic wall, the axilla, and the neck. Breast. The breast consists of mammary glands and associated skin and connective tissues. The mammary glands are modified sweat glands in the superficial fascia anterior to the pectoral muscles and the anterior thoracic wall, figure 3.16. The mammary glands consist of a series of ducts and associated secretory lobules. These converge to form 15 to 20 lactiferous ducts, which open independently onto the nipple. The nipple is surrounded by a circular pigmented area of skin termed the areola. A well-developed connective tissue stroma surrounds the ducts and lobules of the mammary gland. In certain regions, this condenses to form well-defined ligaments, the suspensory ligaments of breast, which are continuous with the dermis of the skin and support the breast. Carcinoma of the breast creates tension on these ligaments, causing pitting of the skin. In non-lactating women, the predominant component of the breast is fat, while glandular tissue is more abundant in lactating women. The breast lies on deep fascia related to the pectoralis major muscle and other surrounding muscles. A layer of loose connective tissue, the retromammary space, separates the breast from the deep fascia and provides some degree of movement over underlying structures. The base or attached surface of each breast extends vertically from ribs to vi, and transversely from the sternum to as far laterally as the mid-axillary line. arterial supply. The breast is related to the thoracic wall and to structures associated with the upper limb. Therefore, vascular supply and drainage can occur by multiple routes. Figure 3.16. Laterally, vessels from the axillary artery, superior thoracic, thoracoacromial, lateral thoracic, and subscapular arteries. Medially, branches from the internal thoracic artery and the second to fourth intercostal arteries via branches that perforate the thoracic wall and overlying muscle. Venous drainage. Veins draining the breast parallel the arteries and ultimately drain into the axillary, internal thoracic, and intercostal veins. Innervation. Innervation of the breast is via anterior and lateral cutaneous branches of the second to sixth intercostal nerves. The nipple is innervated by the fourth intercostal nerve. Lymphatic drainage. Lymphatic drainage of the breast is as follows. Approximately 75% is via lymphatic vessels that drain laterally and superiorly into axillary nodes, figure 3.16. Most of the remaining drainage is into peristernal nodes deep to the anterior thoracic wall and associated with the internal thoracic artery. Some drainage may occur via lymphatic vessels that follow the lateral branches of posterior intercostal arteries and connect with intercostal nodes situated near the heads and necks of ribs. Axillary nodes drain into the subclavian trunks, peristernal nodes drain into the bronchomediastinal trunks, and intercostal nodes drain either into the thoracic duct or into the bronchomediastinal trunks. In the clinic, axillary tail of breast. It is important for clinicians to remember when evaluating the breast for pathology that the upper lateral region of the breast can project around the lateral margin of the pectoralis major muscle and into the axilla. This axillary process, axillary tail, may perforate deep fascia and extend as far superiorly as the apex of the axilla. In the clinic, the breast in men is rudimentary and consists only of small ducts, often composed of cords of cells that normally do not extend beyond the areola. Breast cancer can occur in men. Breast cancer is one of the most common malignancies in women. It develops in the cells of the acini lactiferous ducts and lobules of the breast. Tumor growth and spread depends on the exact cellular site of origin of the cancer. These factors affect the response to surgery, chemotherapy, and radiotherapy. Breast tumors spread via the lymphatics and veins, or by direct invasion. When a patient has a lump in the breast, a diagnosis of breast cancer is confirmed by a biopsy and histological evaluation. Once confirmed, the clinician must attempt to stage the tumor. Staging the tumor means defining the size of the primary tumor, breast cancer, in number and sites of lymph node spread, and the exact site of the primary tumor. Computed tomography CT scanning of the body may be carried out to look for any spread to the lungs, pulmonary metastases, liver, hepatic metastases, or bony metastases, organs to which the tumor may have spread. Breast in men. Further imaging may include bone scanning using radioactive isotopes, which are avidly taken up by the tumor. Metastases in bone, and PETCT, which can visualize active foci of the metastatic disease in the body. Lymph drainage of the breast is complex. Lymph vessels pass to axillary, supraclavicular, and peristernal nodes, and may even pass to abdominal lymph nodes as well as to the opposite breast. Containment of nodal metastatic breast cancer is therefore potentially difficult because it can spread through many lymph node groups. Subcutaneous lymphatic obstruction and tumor growth pull on connective tissue ligaments in the breast, resulting in the appearance of an orange peel texture, pod orange, on the surface of the breast. Further subcutaneous spread can induce a rare manifestation of breast cancer that produces a hard, woody texture to the skin, cancer en cuirasse. A mastectomy, surgical removal of the breast, involves excision of breast tissue. Within the axilla, the breast tissue must be removed from the medial axillary wall. Closely applied to the medial axillary wall is the long thoracic nerve. Damage to this nerve can result in paralysis of the serratus anterior muscle, producing a characteristic winged scapula. It is also possible to damage the nerve to the latissimus dorsi muscle, and this may affect extension, medial rotation, and adduction of the humerus, muscles of the pectoral region, pectoralis major. Each pectoral region contains the pectoralis major, pectoralis minor, and subclavius muscles, figure 3.17 and table 3.1. All originate from the anterior thoracic wall and insert into bones of the upper limb. The pectoralis major muscle is the largest and most superficial of the pectoral region muscles. It directly underlies the breast and is separated from it by deep fascia and the loose connective tissue of the retromammary space. Table 3.1, muscle, pectoralis, major subclavius pectoralis, minor muscles of the pectoral region origin, medial half of clavicle and anterior surface of sternum, first 7 costal cartilages, aponeurosis of external oblique rib eye at junction between rib and costal cartilage, anterior surfaces of the 3rd, 4th, and 5th ribs, and deep fascia overlying the related intercostal spaces, insertion lateral, lip of intertubercular sulcus of humerus, groove on inferior surface of middle third of clavicle coracoid, process of scapula innervation, medial and lateral pectoral nerves, nerve to subclavius medial pectoral nerves, function adduction. Medial rotation and flexion of the humerus at the shoulder joint pulls clavicle medially to stabilize sternoclavicular joint. Depresses tip of shoulder, protracts scapula. The pectoralis major has a broad origin that includes the anterior surfaces of the medial half of the clavicle, the sternum, and related costal cartilages. The muscle fibers converge to form a flat tendon, which inserts into the lateral lip of the intertubercular sulcus of the humerus. The pectoralis major adducts, flexes, and medially rotates the arm, subclavius and pectoralis minor muscles. The subclavius and pectoralis minor muscles underlie the pectoralis major. The subclavius is small and passes laterally from the anterior and medial part of rib to the inferior surface of the clavicle. The pectoralis minor passes from the anterior surfaces of ribs to 2nd to V to the coracoid process of the scapula. Both the subclavius and pectoralis minor pull the tip of the shoulder inferiorly. A continuous layer of deep fascia, the clavipectoral fascia, encloses the subclavius and pectoralis minor and attaches to the clavicle above and to the floor of the axilla below. The muscles of the pectoral region form the anterior wall of the axilla, a region between the upper limb and the neck through which all major structures pass. Nerves, vessels, and lymphatics that pass between the pectoral region and the axilla pass through the clavipectoral. Fascia between the subclavius and pectoralis minor, or pass under the inferior margins of the pectoralis major and minor. Thoracic wall. The thoracic wall is segmental in design and composed of skeletal elements and muscles. It extends between the superior thoracic aperture, bordered by vertebra T ribos in the manubrium of the sternum, and the inferior thoracic aperture, bordered by vertebra TXII, rib swells, the end of rib sheath, the costal margin, and the xiphoid process of the sternum. Skeletal framework. The skeletal elements of the thoracic wall consist of the thoracic vertebrae, intervertebral discs, ribs, and sternum. Thoracic vertebrae. There are 12 thoracic vertebrae, each of which is characterized by articulations with ribs. Typical thoracic vertebra. A typical thoracic vertebra has a heart-shaped vertebral body with roughly equal dimensions in the transverse and anteroposterior directions and a long spinous process, figure 3.18. The vertebral foramen is generally circular, and the laminae are broad and overlap with those of the vertebra below. The superior articular processes are flat, with their articular surfaces facing almost directly posteriorly, while the inferior articular processes project from the laminae and their articular facets face anteriorly. The transverse processes are club-shaped and project posterolaterally. Articulation with ribs. A typical thoracic vertebra has 3 sites on each side for articulation with ribs. 2 demifacets, i.e. partial facets, are located on the superior and inferior aspects of the body for articulation with corresponding sites on the heads of adjacent ribs. The superior costal facet articulates with part of the head of its own rib, and the inferior costal facet articulates with part of the head of the rib below. An oval facet, transverse costal facet, at the end of the transverse process, articulates with the tubercle of its own rib. Not all vertebrae articulate with ribs in the same fashion. Figure 3.19, the superior costal facets on the body of vertebra Ti are complete and articulate with a single facet on the head of its own rib. In other words, the head of rib I does not articulate with vertebra Cvi. Similarly, vertebra Tx and often Tix articulates only with its own ribs and therefore lacks inferior demifacets on the body and vertebrae. Txi and Txii articulate only with the heads of their own ribs. They lack transverse costal facets and have only a single complete facet on each side of their bodies, ribs. There are 12 pairs of ribs, each terminating anteriorly in a costal cartilage, figure 3.20. Although all ribs articulate with the vertebral column, only the costal cartilages of the upper 7 ribs, known as true ribs, articulate directly with the sternum. The remaining 5 pairs of ribs are false ribs. The costal cartilages of rib 7 to X articulate anteriorly with the costal cartilages of the ribs above, and ribs C and Chul have no anterior connection with other ribs or with the sternum and are often called floating ribs. A typical rib consists of a curved shaft with anterior and posterior ends, figure 3.21. The anterior end is continuous with its costal cartilage. The posterior end articulates with the vertebral column and is characterized by a head, neck, and tubercle. Fig. 3.1. 9 atypical thoracic vertebrae. Figure 3.2. 1 a typical rib. A. Anterior view. B. Posterior view of proximal end of rib. The head is somewhat expanded and typically presents 2 articular surfaces separated by a crest. The smaller superior surface articulates with the inferior costal facet on the body of the vertebra above, whereas the larger inferior facet articulates with the superior costal facet of its own vertebra. The neck is a short, flat region of bone that separates the head from the tubercle. The tubercle projects posteriorly from the junction of the neck with the shaft and consists of 2 regions, an articular part and a non-articular part. The articular part is medial and has an oval facet for articulation with a corresponding facet on the transverse process of the associated vertebra. The raised non-articular part is roughened by ligament attachments, scalene tubercle, head-neck tubercle, grooves. The shaft is generally thin and flat with internal and external surfaces. The superior margin is smooth and rounded, whereas the inferior margin is sharp. The shaft bends forward just laterally to tubercle at a site termed the angle. It also has a gentle twist around its longitudinal axis, so that the external surface of the anterior part of the shaft faces somewhat superiorly relative to the posterior part. The inferior margin of the internal surface is marked by a distinct costal groove. Distinct features of upper and lower ribs. The upper and lower ribs have distinct features. Figure 3.22, ribeye. Ribeye is flat in the horizontal plane and has broad superior and inferior surfaces. From its articulation with vertebra Ti, it slopes inferiorly to its attachment to the manubrium of the sternum. The head articulates only with the body of vertebra Ti and therefore has only 1 articular surface. Like other ribs, the tubercle has a facet for articulation with the transverse process. The superior surface of the rib is characterized by a distinct tubercle, the scalene tubercle, which separates 2 smooth grooves that cross the rib approximately midway along the shaft. The anterior groove is caused by the subclavian vein, and the posterior groove is caused by the subclavian artery. Anterior and posterior are Ib12 costal cartilage. Fig. 3.2, 2 atypical ribs. To these grooves, the shaft is roughened by muscle and ligament attachments. Rib 2, like rib or, is flat but twice as long. It articulates with the vertebral column in a way typical of most ribs. Rib 10th, the head of rib X, has a single facet for articulation with its own vertebra. Ribs C and 12th, ribs C and articulate only with the bodies of their own vertebrae and have no tubercles or necks. Both ribs are short, have little curve, and are pointed anteriorly. Sternum. The adult sternum consists of three major elements: the broad and superiorly positioned manubrium of the sternum, the narrow and longitudinally oriented body of the sternum, and the small and inferiorly positioned xiphoid process, figure 3.23, manubrium of the sternum. The manubrium of the sternum forms part of the bony framework of the neck and the thorax. The superior surface of the manubrium is expanded laterally and bears a distinct and palpable notch, the jugular notch, suprasternal notch, in the midline. On either side of this notch is a large oval fossa for articulation with the clavicle. Immediately inferior to this fossa, on each lateral surface of the manubrium, is a facet for the attachment of the first costal cartilage. At the lower end of the lateral border is a demifacet for articulation with the upper half of the interior end of the second costal cartilage, body of the sternum. The body of the sternum is flat. The anterior surface of the body of the sternum is often marked by transverse ridges that represent lines of fusion between the segmental elements called sternobrae, from which this part of the sternum arises embryologically. The lateral margins of the body of the sternum have articular facets for costal cartilages. Superiorly, each lateral margin has a demifacet for articulation with the inferior aspect of the second costal cartilage. Inferior to this demifacet are four facets for articulation with the costal cartilages of ribs 2 to 6. At the inferior end of the body of the sternum is a demifacet for articulation with the upper demifacet on the seventh costal cartilage. The inferior end of the body of the sternum is attached to the xiphoid process. Xiphoid process. The xiphoid process is the smallest part of the sternum. Its shape is variable. It may be wide, thin, pointed, bifid, curved, or perforated. It begins as a cartilaginous structure, which becomes ossified in the adult. On each side of its upper lateral margin is a demifacet for articulation with the inferior end of the seventh costal cartilage, joints, costovertebral joints. A typical rib articulates with and the bodies of adjacent vertebrae, forming a joint with the head of the rib and the transverse process of its related vertebra, forming a costotransverse joint, figure 3.24. Together, the costovertebral joints and related ligaments allow the necks of the ribs either to rotate around their longitudinal axis, which occurs mainly in the upper ribs, or to ascend and descend relative to the vertebral column, which occurs mainly in the lower ribs. The combined movements of all of the ribs on the vertebral column are essential for altering the volume of the thoracic cavity during breathing. Joint with head of rib, the two facets on the head of the rib articulate with the superior facet on the body of its own vertebra, and with the inferior facet on the body of the vertebra above. This joint is divided into two synovial compartments by an intra-articular ligament, which attaches the crest to the adjacent intervertebral disc and separates the two articular surfaces on the head of the rib. The two synovial compartments and the intervening ligament are surrounded by a single joint. Figure 3.2, four costovertebral joints. Capsule attached to the outer margins of the combined articular surfaces of the head and vertebral column. Costotransverse joints. Costotransverse joints are synovial joints between the tubercle of a rib and the transverse process of the related vertebra, figure 3.24. The capsule surrounding each joint is thin. The joint is stabilized by two strong extracapsular ligaments that span the space between the transverse process and the rib on the medial and lateral sides of the joint. The costotransverse ligament is medial to the joint and attaches the neck of the rib to the transverse process. The lateral costotransverse ligament is lateral to the joint and attaches the tip of the transverse process to the rough and non-articular part of the tubercle of the rib. A third ligament, the superior costotransverse ligament, attaches the superior surface of the neck of the rib to the transverse process of the vertebra above. Slight gliding movements occur at the costotransverse joints, sternocostal joints. The sternocostal joints are joints between the upper 7 costal cartilages and the sternum, figure 3.25. The joint between ribway and the manubrium is not synovial and consists of a fibrocartilaginous connection between the manubrium and the costal cartilage. The 2nd to 7th joints are synovial and have thin capsules reinforced by surrounding sternocostal ligaments. The joint between the 2nd costal cartilage and the sternum is divided into 2 compartments by an intra-articular ligament. This ligament attaches the 2nd costal cartilage to the junction of the manubrium and the body of the sternum. Interchondral joints. Interchondral joints occur between the costal cartilages of adjacent ribs, figure 3.25, mainly between the costal cartilages of ribs 7 to X, but may also involve the costal cartilages of ribs V and 6th. Interchondral joints provide indirect anchorage to the sternum and contribute to the formation of a smooth inferior costal margin. They are usually synovial, and the thin fibrous capsules are reinforced by interchondral ligaments. Manubriosternal and xiphisternal joints. The joints between the manubrium and the body of the sternum, and between the body of the sternum and the xiphoid process, are usually symphyses figure 3.25. Only slight angular movements occur between the manubrium and the body of the sternum during respiration. The joint between the body of the sternum and the xiphoid process often becomes ossified with age. A clinically useful feature of the manubriosternal joint is that it can be palpated easily. This is because the manubrium normally angles posteriorly on the body of the sternum, forming a raised feature referred to as the sternal angle. This elevation marks the site of articulation of rib 2 with the sternum. Rib I is not palpable because it lies inferior to the clavicle and is embedded in tissues at the base of the neck. Therefore, rib 2 is used as a reference for counting ribs and can be felt immediately lateral to the sternal angle. In addition, the sternal angle lies on a horizontal plane that passes through the intervertebral disc between vertebrae TIV and TV, see figure 3.10. This plane separates the superior mediastinum from the inferior mediastinum and marks the superior border of the pericardium. The plane also passes through the end of the ascending aorta, and the beginning of the arch of the aorta, the end of the arch of the aorta, and the beginning of the thoracic aorta, and the bifurcation of the trachea, and just superior to the pulmonary trunk. See figure 3.79 and 3.86. Intercostal spaces. Intercostal spaces lie between adjacent ribs and are filled by intercostal muscles, figure 3.26. Intercostal nerves and associated major arteries and veins lie in the costal groove along the inferior margin of the superior rib and pass in the plane between the inner 2 layers of muscles. In each space, the vein is the most superior structure and is therefore highest in the costal groove. The artery is inferior to the vein, and the nerve is inferior to the artery and often not protected by the groove. Therefore, the nerve is the structure most at risk when objects perforate the upper aspect of an intercostal space. Small collateral branches of the major intercostal nerves and vessels are often present superior to the inferior rib below, deep to the intercostal spaces and ribs, and separating these structures from the underlying pleura is a layer of loose connective tissue called endothoracic fascia, which contains variable amounts of fat. Superficial to the spaces are deep fascia, superficial fascia, and skin. Muscles associated with the upper limbs and back overlie the spaces. In the clinic, cervical ribs. Cervical ribs are present in approximately 1% of the population. A cervical rib is an accessory rib articulating with vertebra CVII. The anterior end attaches to the superior border of the anterior aspect of rib I. Plain radiographs may demonstrate cervical ribs as small horn-like structures. See Figure 3.106. It is often not appreciated by clinicians that a fibrous band commonly extends from the anterior tip of the small cervical ribs to rib eye, producing a cervical band that is not visualized on radiography. In patients with cervical ribs and cervical bands, structures that normally pass over rib eye, see Figure 3.7, are elevated by and pass over the cervical rib and band. Clinically, thoracic outlet syndrome is used to describe symptoms resulting from abnormal compression of the brachial plexus of nerves as it passes over the first rib and through the axillary inlet into the upper limb. The anterior ramus of T1 passes superiorly out of the superior thoracic aperture to join and become part of the brachial plexus. Cervical band from a cervical rib is one cause of thoracic outlet syndrome by putting upward stresses on the lower parts of the brachial plexus as they pass over the cervical band and related cervical rib. Fig. 3.26 intercostal space. A. Anterolateral view. B. Details of an intercostal space and relationships. In the clinic, collection of sternal bone marrow. The subcutaneous position of the sternum makes it possible to place a needle through the hard outer cortex into the internal or medullary cavity containing bone marrow. Once the needle is in this position, bone marrow can be aspirated. Evaluation of this material under the microscope helps clinicians diagnose certain blood diseases such as leukemia. In the clinic, rib fractures. Single rib fractures are of little consequence, though extremely painful. After severe trauma, ribs may be broken in 2 or more places. If enough ribs are broken, a loose segment of chest wall, a flail segment, flail chest, is produced. When the patient takes a deep inspiration, the flail segment moves in the opposite direction to the chest wall, preventing full lung expansion and creating a paradoxically moving segment. If a large enough segment of chest wall is affected, ventilation may be impaired and assisted ventilation may be required until the ribs have healed. Muscles of the thoracic wall include those that fill and support the intercostal spaces, those that pass between the sternum and the ribs, and those that cross several ribs between costal attachments. Table 3.2. The muscles of the thoracic wall, together with muscles between the vertebrae and ribs posteriorly, i.e. the levator costarum and serratus posterior superior and serratus posterior inferior muscles, alter the position of the ribs and sternum, and so change the thoracic volume during breathing. They also reinforce the thoracic wall. Intercostal muscles. The intercostal muscles are 3 flat muscles found in each intercostal space that pass between adjacent ribs, Figure 3.27. Individual muscles in this group are named according to their positions. When external intercostal muscles are the most superficial. The internal intercostal muscles are sandwiched between the external and innermost muscles. The innermost intercostal muscles are the deepest of the 3 muscles. Thorax. Table 3.2. Muscles of the thoracic wall muscle. External intercostal, internal intercostal, innermost intercostal, subcostales, transversus. Thoracic superior attachment, inferior margin of rib above lateral edge of costal groove of rib above medial edge of costal groove of rib above internal surface near angle. Of lower ribs, inferior margins, internal surfaces of costal cartilages of 2nd to 6th ribs, inferior attachment, superior margin of rib below. Superior margin of rib below deep to the attachment of the related external intercostal internal aspect of superior margin of rib below internal surface of 2nd or 3rd rib below inferior aspect of deep surface of body of sternum, xiphoid process, and costal cartilages of ribs of innervation, intercostal nerves, T1, T11 intercostal nerves, T1, T11 intercostal nerves, T1, T11 related intercostal nerves function most active during inspiration, supports intercostal space, moves ribs superiorly, most active during expiration, supports intercostal space, Moves ribs inferiorly, acts with internal intercostal muscles, may depress ribs, depresses costal cartilages. The intercostal muscles are innervated by the related intercostal nerves. As a group, the intercostal muscles provide structural support for the intercostal spaces during breathing. They can also move the ribs. External intercostal muscles. The 11 pairs of external intercostal muscles extend from the inferior margins, lateral edges of costal grooves of the ribs above, to the superior margins of the ribs below. When the thoracic wall is viewed from a lateral position, the muscle fibers pass obliquely anteroinferiorly, figure 3.27. The muscles extend around the thoracic wall from the regions of the tubercles of the ribs to the costal cartilages, where each layer continues as a thin connective tissue, aponeurosis, termed the external intercostal membrane. The external intercostal muscles are most active in inspiration. Internal intercostal muscles. The 11 pairs of internal intercostal muscles pass between the most inferior lateral edge of the costal grooves of the ribs above to the superior margins of the ribs below. They extend from parasternal regions where the muscles course between adjacent costal cartilages to the angle of the ribs posteriorly, figure 3.27. This layer continues medially toward the vertebral column in each intercostal space as the internal intercostal membrane. The muscle fibers pass in the opposite direction to those of the external intercostal muscles. When the thoracic wall is viewed from a lateral position, the muscle fibers pass obliquely posterior-inferiorly. The internal intercostal muscles are most active during expiration. Innermost intercostal muscles. The innermost intercostal muscles are the least distinct of the intercostal muscles, and the fibers have the same orientation as the internal intercostals, figure 3.27. These muscles are most evident in the lateral thoracic wall. They extend between the inner surfaces of adjacent ribs, from the medial edge of the costal groove to the deep surface of the rib below. Importantly, the neurovascular bundles associated with the intercostal spaces pass around the thoracic wall and the costal grooves in a plane between the innermost and internal intercostal muscles, subcostales. The subcostales are in the same plane as the innermost intercostals, span multiple ribs, and are more numerous in lower regions of the posterior thoracic wall, figure 3.28a. They extend from the internal surfaces of one rib to the internal surface of the second, next or third rib below. Their fibers parallel the course of the internal intercostal, fig 3.28a subcostal muscles, b transversus thoracis muscles, and extend from the angle of the ribs to more medial positions on the ribs below. Transversus thoracis muscles. The transversus thoracis muscles are found on the deep surface of the anterior thoracic wall, figure 3.28b, and in the same plane as the innermost intercostals. The transversus thoracis muscles originate from the posterior aspect of the xiphoid process, the inferior part of the body of the sternum, and the adjacent costal cartilages of the lower true ribs. They pass superiorly and laterally to insert into the lower borders of the costal cartilages of ribs 2 to 6. They most likely pull these latter elements inferiorly. The transversus thoracis muscles lie deep to the internal thoracic vessels and secure these vessels to the wall. Arterial supply. Vessels that supply the thoracic wall consist mainly of posterior and anterior intercostal arteries, which pass around the wall between adjacent ribs and intercostal spaces, figure 3.29. These arteries originate from the aorta and internal thoracic arteries, which in turn arise from the subclavian arteries in the root of the neck. Together, the intercostal arteries form a basket-like pattern of vascular supply around the thoracic wall. Posterior intercostal arteries. Posterior intercostal arteries originate from vessels associated with the posterior thoracic wall. The upper two posterior intercostal arteries on each side are derived from the supreme intercostal artery, which descends into the thorax as a branch of the costocervical trunk in the neck. The costocervical trunk is a posterior branch of the subclavian artery, figure 3.29. 156 figure 3.29 arteries of the thoracic wall. The remaining 9 pairs of posterior intercostal arteries arise from the posterior surface of the thoracic aorta. Because the aorta is on the left side of the vertebral column, those posterior intercostal vessels passing to the right side of the thoracic wall cross the midline anterior to the bodies of the vertebrae, and therefore are longer than the corresponding vessels on the left. In addition to having numerous branches that supply various components of the wall, the posterior intercostal arteries have branches that accompany lateral cutaneous branches of the intercostal nerves to superficial regions, anterior intercostal arteries. The anterior intercostal arteries originate directly or indirectly as lateral branches from the internal thoracic arteries. Figure 3.29. Each internal thoracic artery arises as a major branch of the subclavian artery in the neck. It passes anteriorly over the cervical dome of the pleura and descends vertically through the superior thoracic aperture and along the deep aspect of the anterior thoracic wall. On each side, the internal thoracic artery lies posterior to the costal cartilages of the upper 6 ribs and about 1 centimeter lateral to the sternum. At approximately the level of the 6th intercostal space, it divides into 2 terminal branches: the superior epigastric artery, which continues inferiorly into the anterior abdominal wall, figure 3.29, and the musculophrenic artery, which passes along the costal margin, goes through the diaphragm, and ends near the last intercostal space. Anterior intercostal arteries that supply the upper 6 intercostal spaces arise as lateral branches from the internal thoracic artery, whereas those supplying the lower spaces arise from the musculophrenic artery. In each intercostal space, the anterior intercostal arteries usually have 2 branches. One passes below the margin of the upper rib. The other passes above the margin of the lower rib and meets a collateral branch of the posterior intercostal artery. The distributions of the anterior and posterior intercostal vessels overlap and can develop anastomotic connections. The anterior intercostal arteries are generally smaller than the posterior vessels. In addition to anterior intercostal arteries and a number of other branches, the internal thoracic arteries give rise to perforating branches that pass directly forward between the costal cartilages to supply structures external to the thoracic wall. These vessels travel with the anterior cutaneous branches of the intercostal nerves. Venous drainage. Venous drainage from the thoracic wall generally parallels the pattern of arterial supply, figure 3.30. Centrally, the intercostal veins ultimately drain into the zygous system of veins or into internal thoracic veins, which connect with the brachiocephalic veins in the neck. Often the upper posterior intercostal veins on the left side come together and form the left superior intercostal vein, which empties into the left brachiocephalic vein. Similarly, the upper posterior intercostal veins on the right side may come together and form the right superior intercostal vein, which empties into the azygos vein. Lymphatic drainage. Lymphatic vessels of the thoracic wall drain mainly into lymph nodes associated with the internal thoracic arteries' peristernal nodes, with heads and necks of ribs, intercostal nodes, and with the diaphragmatic nodes, figure 3.31. Diaphragmatic nodes are posterior to the xiphoid and at sites where the phrenic nerves penetrate the diaphragm. They also occur in regions where the diaphragm is attached to the vertebral column. Peristernal nodes drain into bronchomediastinal trunks. Intercostal nodes in the upper thorax also drain into bronchomediastinal trunks, whereas intercostal nodes in the lower thorax drain into the thoracic duct. Nodes associated with the diaphragm interconnect with peristernal, prevertebral, and juxtaesophageal nodes, brachiocephalic nodes, anterior to the brachiocephalic veins in the superior mediastinum, and lateral aortic lumbar nodes in the abdomen. Superficial regions of the thoracic wall drain mainly into axillary lymph nodes in the axilla or peristernal nodes. Innervation intercostal nerves. Innervation of the thoracic wall is mainly by the intercostal nerves, which are the anterior rami of spinal nerves, T1 to T11, and lie in the intercostal spaces between adjacent ribs. The anterior ramus of spinal nerve, T12, subcostal nerve, is inferior to rib 5, figure 3.32. A typical intercostal nerve passes laterally around the thoracic wall in an intercostal space. The largest of the branches is the lateral cutaneous branch, which pierces the lateral thoracic wall and divides into an anterior branch and a posterior branch that innervate the overlying skin. The intercostal nerves end as anterior cutaneous branches, which emerge either peristernally between adjacent costal cartilages or laterally to the midline on the anterior abdominal wall to supply the skin. In addition to these major branches, small collateral branches can be found in the intercostal space running along the superior border of the lower rib. In the thorax, the intercostal nerves carry somatic motor innervation to the muscles of the thoracic wall, intercostal, subcostal, and transversus thoracis muscles, somatic sensory innervation from the skin and parietal pleura, and postganglionic sympathetic fibers to the periphery. Figure 3.32, intercostal nerves. Sensory innervation of the skin overlying the upper thoracic wall is supplied by cutaneous branches, supraclavicular nerves, which descend from the cervical plexus in the neck. In addition to innervating the thoracic wall, intercostal nerves innervate other regions. The anterior ramus of T1 contributes to the brachial plexus. In the clinic, surgical access to the chest. A surgical access is potentially more challenging in the chest given the rigid nature of the thoracic cage. Moreover, access is also dependent upon the organ that is operated upon and its relationships to subdiaphragmatic structures and structures in the neck. The most common approaches are a median sternotomy and a lateral thoracotomy. A median sternotomy involves making a vertical incision in the sternum from just below the sternal notch to the distal end of the xiphoid process. Care must be taken not to cause injury to the vessels, in particular to the brachiocephalic veins. Bleeding from the branches of the internal thoracic artery can occur and needs to be controlled. Opening the sternum causes traction on the upper ribs and may lead to rib fractures. Sometimes partial sternotomy is performed. The lateral cutaneous branch of the second intercostal nerve, the intercostal brachial nerve, contributes to cutaneous innervation of the medial surface of the upper arm. The lower intercostal nerves supply the muscles, skin, and peritoneum of the abdominal wall, with the incision involving only the upper part of the sternum and ending at the level of manubriosternal junction or just below. A median sternotomy allows access to the heart, including coronary arteries and valves, pericardium, great vessels, anterior mediastinum, and thymus, as well as to the lower trachea. It can also be used for removal of retrosternal goiter or during esophagectomy. The incision can be extended laterally into the supraclavicular region, giving access to the subclavian and carotid arteries. A lateral thoracotomy gives access to the ipsilateral hemithorax and its contents, including the lung, mediastinum, esophagus, and heart. Left lateral thoracotomy, figure 3.33. However, it involves division of muscles of the thoracic wall, which leads to significant postoperative pain that needs to be well controlled to avoid restricted lung function. The figure 3.3. 3 right thoracotomy for esophageal cancer with intrathoracic large bore drain. In this case, a neoesophagus has been fashioned from the stomach. Continues. In the clinic, Kant. Incision starts at the anterior axillary line and then passes below the tip of the scapula and is extended superiorly between the posterior midline and medial border of the scapula. The pleural cavity is entered through an intercostal space. In older patients and those with osteoporosis, a short segment of rib is often resected to minimize the risk of a rib fracture. In the clinic, thoracostomy chest tube insertion. Insertion of a chest tube is a commonly performed procedure and is indicated to relieve air or fluid trapped in the thorax between the lung and the chest wall pleural cavity. This procedure is done for pneumothorax, hemopneumothorax, malignant pleural effusion emphysema, hydrothorax, and chylothorax, and also after thoracic surgery. Chest tube insertion is now commonly done with direct ultrasound guidance. This approach allows the physician both to assess whether the pleural effusion is simple or complex and loculated, and to select the safest site for entering the pleural space. In some cases of pneumothorax, a chest drain can be inserted under computed tomography guidance, especially in patients with underlying lung disease where it is difficult to differentiate a large bulla from free air in the pleural space. The position of the thoracostomy tube is usually between the anterior axillary and mid-axillary anatomical lines from anterior to posterior, and in either the fourth or fifth intercostal space. The position of the ribs in this region should be clearly marked. Anesthetic should be applied to the superior border of the rib and the inferior aspect of the intercostal space, including one ribbon space above and one ribbon space below. The neurovascular bundle runs in the neurovascular plane, which lies in the superior aspect of the intercostal space just below the rib. Hence, the reason for positioning the tube on the superior border of a rib, i.e. at the lowest position in the intercostal space. Minimally invasive thoracic surgery, video-assisted thoracic surgery VATS, involves making small 1 cm incisions in the intercostal spaces, placing a small camera on a telescope, and manipulating other instruments through additional small incisions. A number of procedures can be performed in this manner, including lobectomy, lung biopsy, and esophagectomy in the clinic. Intercostal nerve block. Local anesthesia of intercostal nerves produces excellent analgesia in patients with chest trauma, and in those patients requiring anesthesia for a thoracotomy, mastectomy, or upper abdominal surgical procedures. The intercostal nerves are situated inferior to the rib borders in the neurovascular bundle. Each neurovascular bundle is situated deep to the external and internal intercostal muscle groups. The nerve block may be undertaken using a blind technique or under direct imaging guidance. The patient is placed in the appropriate position to access the rib. Typically, under ultrasound guidance, a needle may be advanced into the region of the subcostal groove, followed by an injection with a local anesthetic. Depending on the type of anesthetic used, analgesia may be short or long-acting. Given the position of the neurovascular bundle and the subcostal groove, complications may include puncture of the parietal pleura and an ensuing pneumothorax. Bleeding may also occur if the artery or vein is damaged during the procedure. Diaphragm. The diaphragm is a thin musculotendinous structure that fills the inferior thoracic aperture and separates the thoracic cavity from the abdominal cavity, figure 3.34 and see chapter 4. It is attached peripherally to the xiphoid process of the sternum, costal margin of the thoracic wall, and ends of ribs Shi and Shu, ulna ligaments that span across structures of the posterior abdominal wall and vertebrae of the lumbar region. From these peripheral attachments, muscle fibers converge to join the central tendon. The pericardium is attached to the middle part of the central tendon. In the median sagittal plane, the diaphragm slopes inferiorly from its anterior attachment to the xiphoid, approximately at vertebral level, TVII, to its posterior attachment to median arcuate ligament, crossing anteriorly to the aorta at approximately vertebral level, TXII. Structures traveling between the thorax and abdomen pass through the diaphragm or between the diaphragm and its peripheral attachments. The inferior vena cava passes through the central tendon at approximately vertebral level, TVII. Figure 3.34 diaphragm. Thorax. An esophagus passes through the muscular part of the diaphragm, just to the left of midline, approximately at vertebral level, TX. The vagus nerves pass through the diaphragm with the esophagus. The aorta passes behind The posterior attachment of the diaphragm at vertebral level, TXII. The thoracic duct passes behind the diaphragm with the aorta. The azygos and hemiazygos veins may also pass through the aortic hiatus or through the crura of the diaphragm. Other structures outside the posterior attachments of the diaphragm lateral to the aortic hiatus include the sympathetic trunks. The greater, lesser, and least splanchnic nerves penetrate the crura. Arterial supply. The arterial supply to the diaphragm is from vessels that arise superiorly and inferiorly to it. See figure 3.34. From above, pericardicophrenic and musculophrenic arteries supply the diaphragm. These vessels are branches of the internal thoracic arteries. Superior phrenic arteries, which arise directly from lower parts of the thoracic aorta, and small branches from intercostal arteries contribute to the supply. The largest arteries supplying the diaphragm arise from below it. These arteries are the inferior phrenic arteries, which branch directly from the abdominal aorta. Venous drainage. Venous drainage of the diaphragm is by veins that generally parallel the arteries. The veins drain into the brachiocephalic veins in the neck, the azygos system of veins, or content abdominal veins, left suprarenal vein, and inferior vena cava. Innervation. The diaphragm is innervated by the phrenic nerves C3, C4, and C5, which penetrate the diaphragm and innervated from its abdominal surface. Contraction of the domes of the diaphragm flattens the diaphragm, thereby increasing thoracic volume. Movements of the diaphragm are essential for normal breathing. Movements of the thoracic wall and diaphragm during breathing. One of the principal functions of the thoracic wall and the diaphragm is to alter the volume of the thorax and thereby move air in and out of the lungs. During breathing, the dimensions of the thorax change in the vertical, lateral, and anteroposterior directions. Elevation and depression of the diaphragm significantly alter the vertical dimensions of the thorax. Depression results when the muscle fibers of the diaphragm contract. Elevation occurs when the diaphragm relaxes. Changes in the anteroposterior and lateral dimensions result from elevation and depression of the ribs. Figure 3.35. The posterior ends of the ribs articulate with the vertebral column, whereas the anterior ends of most ribs articulate with the sternum or adjacent ribs. Because the anterior ends of the ribs are inferior to the posterior ends, when the ribs are elevated, they move the sternum upward and forward. Also, the angle between the body of the sternum and the manubrium may become slightly less acute. When the ribs are depressed, the sternum moves downward and backward. This pump handle movement changes the dimensions of the thorax in the anteroposterior direction, figure 3.35a, as well as the anterior ends of the ribs being lower than the posterior ends. The middles of the shafts tend to be lower than the two ends. When the shafts are elevated, the middles of the shafts move laterally. This bucket handle movement increases the lateral dimensions of the thorax, figure 3.35b. Any muscles attaching to the ribs can potentially move one rib relative to another and therefore act as accessory respiratory muscles. Muscles in the neck and the abdomen can fix or alter the positions of upper and lower ribs. Figure 3.35 movement of thoracic wall during breathing. A. Pump handle movement of ribs and sternum. B. Bucket handle movement of ribs. In the clinic, diaphragmatic paralysis. In cases of phrenic nerve palsy, diaphragmatic paralysis ensues, which is manifested by the elevation of the diaphragm muscle on the affected side, figure 3.36. The most important cause of the phrenic nerve palsy that should never be overlooked is malignant infiltration of the nerve by lung cancer. Other causes include post-viral neuropathy, in particular related to varicella-zoster virus, trauma, iatrogenic injury during thoracic, surgery, and degenerative changes in the cervical spine with compression of the C3-C5 nerve roots. Most patients with unilateral diaphragmatic paralysis are asymptomatic and require no treatment. Some may report shortness of breath, particularly on exertion. Bilateral paralysis of the diaphragm is rare but can cause significant respiratory distress. Surgical plication of the diaphragm can be performed in cases with respiratory compromise and is often done laparoscopically. The surgeon creates folds in the paralyzed diaphragm and sutures them in place, reducing the mobility of the diaphragmatic muscle. There is usually good improvement in lung function, exercise tolerance, and shortness of breath after the procedure. Figure 3.36 chest radiograph, showing an elevated right hemodiaphragm in a patient with right-sided diaphragmatic paralysis, pleural cavities, 2 pleural cavities, one on either side of the mediastinum, surround the lungs, figure 3.37, and superiorly they extend above ribeye into the root of the neck. Inferiorly they extend to a level just above the costal margin. The medial wall of each pleural cavity is the mediastinum pleura. Each pleural cavity is lined by a single layer of flat cells, mesothelium, and an associated layer of supporting connective tissue. Together, they form the pleura. The pleura is divided into 2 major types based on location. Pleura associated with the walls of a pleural cavity is parietal pleura, figure 3.37. Pleura that reflects from the medial wall and onto the surface of the lung is visceral pleura, figure 3.37, which adheres to and covers the lung. Each pleural cavity is the potential space enclosed between the visceral and parietal pleurae. They normally contain only a very thin layer of serous fluid. As a result, the surface of the lung, which is covered by visceral pleura, directly opposes and freely slides over the parietal pleura attached to the wall. Parietal pleura. The names given to the parietal pleura correspond to the parts of the wall with which they are associated. Figure 3.38. Round pleura, related to the ribs and intercostal spaces, is termed the costal part. And pleura covering the diaphragm is the diaphragmatic part, and pleura covering the mediastinum is the mediastinal part. The dome-shaped layer of parietal pleura lining the cervical extension of the pleural cavity is cervical pleura, domopleura, or pleural cupola. Covering the superior surface of the cervical pleura is a distinct dome-like layer of fascia, the suprapleural membrane, figure 3.38. This connective tissue membrane is attached laterally to the medial margin of the first rib and behind to the transverse process of vertebrae vi. Superiorly, the membrane receives muscle fibers from some of the deep muscles in the neck scalene muscles that function to keep the membrane taut. The suprapleural membrane provides apical support for the pleural cavity in the root of the neck. In the region of vertebrae TV to TVII, the mediastinal pleura reflects off the mediastinum as a tubular sleeve-like covering for structures, i.e. airway, vessels, nerves, lymphatics, that pass between the lung and mediastinum. This sleeve-like covering and the structures it contains forms the root of the lung. The root joins the medial surface of the lung at an area referred to as the hilum of the lung. Here, the mediastinal pleura is continuous with the visceral pleura. The parietal pleural is innervated by somatic afferent fibers. The costal pleura is innervated by branches from the intercostal nerves, and pain would be felt in relation to the thoracic wall. The diaphragmatic pleura and the mediastinal pleura are innervated mainly by the phrenic nerves, originating at spinal cord levels C3, C4, and C5. Pain from these areas would refer to the C3, C4, and C5 dermatomes lateral neck and the supraclavicular region of the shoulder. Peripheral reflections. The peripheral reflections of parietal pleura mark the extent of the pleural cavities, figure 3.39. Superiorly, the pleural cavity can project as much as 3 to 4 centimeters above the first costal cartilage, but does not extend above the neck of rib bore. This limitation is caused by the inferior slope of rib bore to its articulation with the manubrium. Anteriorly, the pleural cavities approach each other posterior to the upper part of the sternum. However, posterior to the lower part of the sternum, the parietal pleura does not come as close to the midline on the left side as it does on the right, because the middle mediastinum containing the pericardium and heart bulges to the left. Inferiorly, the costal pleura reflects onto the diaphragm above the costal margin. In the mid-clavicular line, the pleural cavity extends inferiorly to approximately rib 8th. In the mid-axillary line, it extends to rib 10th from this point. The inferior margin courses somewhat horizontally, crossing ribs Xi and Schwoll to reach vertebra Tixii. From the mid-clavicular line to the vertebral column, the inferior boundary of the pleura can be approximated by a line that runs between rib 7, rib X, and vertebra Tixii. Visceral pleura. The visceral pleura is continuous with the parietal pleura at the hilum of each lung, where structures enter and leave the organ. The visceral pleura is firmly attached to the surface of the lung, including both opposed surfaces of the fissures that divide the lungs into lobes. Although the visceral pleura is innervated by visceral afferent nerves that accompany bronchial vessels, pain is generally not elicited from this tissue. Pleural recesses. The lungs do not completely fill the anterior or posterior inferior regions of the pleural cavities, figure 3.40. This results in recesses in which two layers of parietal pleura become opposed. Expansion of the lungs into these spaces usually occurs only during forced inspiration. The recesses also provide potential spaces in which fluids can collect and from which fluids can be aspirated. Costomediastinal recesses. Anteriorly, a costomediastinal recess occurs on each side where costal pleura is opposed to mediastinal pleura. The largest is on the left side in the region overlying the heart, figure 3.40. Costodiaphragmatic recesses. The largest and clinically most important recesses are the costodiaphragmatic recesses, which occur in each pleural cavity between the costal pleura and diaphragmatic pleura, figure 3.40. The costodiaphragmatic recesses are the regions between the inferior margin of the lungs and inferior margin of the pleural cavities. They are deepest after forced expiration and shallowest after forced inspiration. During quiet respiration, the inferior margin of the lung crosses rib 6 in the midclavicular line and rib 7 in the mid-axillary line, and then courses somewhat horizontally to reach the vertebral column at vertebral level TX. Thus, from the midclavicular line and around the thoracic wall to the vertebral column, the inferior margin of the lung can be approximated by a line running between rib 6, rib 7, and vertebra TX. The inferior margin of the pleural cavity at the same points is rib 7, rib X, and vertebra Tixii. The costodiaphragmatic recess is the region between the two margins. During expiration, the inferior margin of the lung rises, and the costodiaphragmatic recess becomes larger. Figure 3.40, parietal pleural reflections and recesses. In the clinic, pleural effusion. A pleural effusion occurs when excess fluid accumulates within the pleural space. As the fluid accumulates within the pleural space, the underlying lung is compromised and may collapse as the volume of fluid increases. Once a pleural effusion has been diagnosed, fluid often will be aspirated to determine the cause, which can include infection, malignancy, cardiac failure, hepatic disease, and pulmonary embolism. A large pleural effusion needs to be drained to allow the collapsed part of the lung to re-expand and improve breathing, figure 3.41. In the clinic, pneumothorax. A pneumothorax is a collection of gas or air within the pleural cavity, figure 3.42. When air enters the pleural cavity, the tissue elasticity of the parenchyma causes the lung to collapse within the chest, impairing the lung function. Occasionally, the gas within the pleural cavity may accumulate to such an extent that the mediastinum is pushed to the opposite side, compromising the other lung. This is termed tension pneumothorax and requires urgent treatment. Most pneumothoraces are spontaneous, i.e. they occur in the absence of no known pathology and no known lung disease. In addition, pneumothoraces may occur as a result of trauma, inflammation, smoking, and other underlying pulmonary diseases. Certain pulmonary metastases, such as in patients with osteosarcoma, may cause spontaneous pneumothorax. especially after chemotherapy. The occurrence of pneumothorax interferes with cancer treatment and increases mortality. The symptoms of pneumothorax are often determined by the degree of air leak and the rate at which the accumulation of gas occurs and the ensuing lung collapses. They include pain, shortness of breath, and cardiorespiratory collapse, if severe. Figure 3.42, pneumothorax in a patient with extensive subcutaneous emphysema, lungs. Two lungs are organs of respiration and lie on either side of the mediastinum, surrounded by the right and left pleural cavities. Air enters and leaves the lungs via main bronchi, which are branches of the trachea. The pulmonary arteries deliver deoxygenated blood to the lungs from the right ventricle of the heart. Oxygenated blood returns to the left atrium via the pulmonary veins. The right lung is normally a little larger than the left lung because the middle mediastinum containing the heart bulges more to the left than to the right. Each lung has a half-cone shape with a base, apex, two surfaces, and three borders, figure 3.43. The base sits on the diaphragm, and the apex projects above rib high and into the root of the neck. With two surfaces, the costal surface lies immediately adjacent to the ribs and intercostal spaces of the thoracic wall. The mediastinal surface lies against the mediastinum anteriorly and the vertebral column posteriorly and contains the comma-shaped hilum of the lung through which structures enter and leave. And the three borders, the inferior border of the lung is sharp and separates the base from the costal surface. The anterior and posterior borders separate the costal surface from the medial surface. Unlike the anterior and inferior borders, which are sharp, the posterior border is smooth and rounded. The lungs lie directly adjacent to and are indented by structures contained in the overlying area. The heart and major vessels form bulges in the mediastinum that indent the medial surfaces of the lung. The ribs indent the costal surfaces. Pathology, such as tumors or abnormalities in one structure, can affect the related structure, root and hilum. The root of each lung is a short tubular collection of structures that together attach the lung to structures in the mediastinum. Figure 3.44. It is covered by a sleeve of mediastinal pleura that reflects onto the surface of the lung as visceral pleura. The region outlined by this pleural reflection on the medial surface of the lung is the hilum, where structures enter and leave. A thin blade-like fold of pleura projects inferiorly from the root of the lung and extends from the hilum to the mediastinum. This structure is the pulmonary ligament. It may stabilize the position of the inferior lobe and may also accommodate the down and up translocation of structures in the root during breathing. In the mediastinum, the vagus nerves pass immediately posterior to the roots of the lungs, while the phrenic nerves pass immediately anterior to them. Within each root and located in the hilum are a pulmonary artery and two pulmonary veins, a main bronchus and bronchial vessels, and nerves and lymphatics. Generally, the pulmonary artery is superior at the hilum, the pulmonary veins are inferior, and the bronchi are somewhat posterior in position. On the right side, the lobar bronchus to the superior lobe branches from the main bronchus in the root, unlike on the left where it branches within the lung itself, and is superior to the pulmonary artery. Right lung. The right lung has three lobes and two fissures, figure 3.45a. Normally, the lobes are freely movable against each other because they are separated almost to the hilum by invaginations of visceral pleura. These invaginations form the fissures. The oblique fissure separates the inferior lobe, lower lobe from the superior lobe and the middle lobe of the right lung. The horizontal fissure separates the superior lobe, upper lobe, from the middle lobe. The approximate position of the oblique fissure on a patient in quiet respiration can be marked by a curved line on the thoracic wall that begins roughly at the spinous process of the vertebrative level of the spine, crosses the fifth interspace laterally, and then follows the contour of rib C anteriorly, CPP 241 to 242, The horizontal fissure follows the fourth intercostal space from the sternum until it meets the oblique fissure as it crosses rib. Fifth, the orientations of the oblique and horizontal fissures determine where clinicians should listen for lung sounds from each lobe. The largest surface of the superior lobe is in contact with the upper part of the anterolateral wall, and the apex of this lobe projects into the root of the neck. The surface of the middle lobe lies mainly adjacent to the lower anterior. Figure 3.4 for roots and hilum of the lungs. 172, figure 3.45a, right lung. B, major structures related to the right lung and lateral wall. The costal surface of the inferior lobe is in contact with the posterior and inferior walls. When listening to lung sounds from each of the lobes, it is important to position the stethoscope on those areas of the thoracic wall related to the underlying positions of the lobe CP243. The medial surface of the right lung lies adjacent to a number of important structures in the mediastinum and the root of the neck, figure 3.45b. These include the heart, inferior vena cava, superior vena cava, azygos vein, and esophagus, the right subclavian artery and vein arch over, and are related to the superior lobe of the right lung as they pass over the dome of the cervical pleura and into the axilla. Left lung. The left lung is smaller than the right lung and has two lobes separated by an oblique fissure, figure 3.46a. The oblique fissure of the left lung is slightly more oblique than the corresponding fissure of the right lung. During quiet respiration, the approximate position of the left oblique fissure can be marked by a curved line on the thoracic wall that begins between the spinous processes of vertebrae Ti and Tiv, crosses the fifth interspace laterally, and follows the contour of rib size anteriorly CPP 241 to 242. As with the right lung, the orientation of the oblique fissure determines where to listen for lung sounds from each lobe. The largest surface of the superior lobe is in contact with the upper part of the anterolateral wall, and the apex of this lobe projects into the root of the neck. The costal surface of the inferior lobe is in contact with the posterior and inferior walls. When listening to lung sounds from each of the lobes, the stethoscope should be placed on those areas of the thoracic wall related to the underlying positions of the lobes CP243. The inferior portion of the medial surface of the left lung, unlike the right lung, is notched because of the heart's projection into the left pleural cavity from the middle mediastinum. From the anterior border of the lower part of the superior lobe, a tongue-like extension, the lingula of the left lung, projects over the heart bulge. The medial surface of the left lung lies adjacent to a number of important structures in the mediastinum and root of the neck, figure 3.46b. These include the heart, aortic arch, thoracic aorta, and esophagus, the left subclavian artery and vein arch over, and are related to the superior lobe of the left lung as they pass over the dome of the cervical pleura and into the axilla. Bronchial tree. The trachea is a flexible tube that extends from vertebral level CVI in the lower neck to vertebral level TIVI in the mediastinum, where it bifurcates into a right and a left main bronchus, figure 3.47. The trachea is held open by C-shaped transverse cartilage rings embedded in its wall, the open part of the C facing posteriorly. The lowest tracheal ring has a hook-shaped structure, the carina, that projects backward in the midline between the origins of the two main bronchi. The posterior wall of the trachea is composed mainly of smooth muscle. Each main bronchus enters the root of a lung and passes through the hilum into the lung itself. The right main bronchus is wider and takes a more vertical course through the root and hilum than the left main bronchus, figure 3.47a. Therefore, inhaled foreign bodies tend to lodge more frequently on the right side than on the left. The main bronchus divides within the lung into lobar bronchi, secondary bronchi, each of which supplies a lobe. On the right side, the lobar bronchus to the superior lobe originates within the root of the lung. The lobar bronchi further divide into segmental bronchi, tertiary bronchi, which supply bronchopulmonary segments, figure 3.47b. Within each bronchopulmonary segment, the segmental bronchi give rise to multiple generations of divisions and ultimately to bronchioles, which further subdivide and supply the respiratory surfaces. The walls of the bronchi are held open by discontinuous, elongated plates of cartilage, but these are not present in bronchioles, bronchopulmonary segments. A bronchopulmonary segment is the area of lung supplied by a segmental bronchus and its accompanying pulmonary artery branch. Tributaries of the pulmonary vein tend to pass intersegmentally between and around the margins of segments. Figure 3.47a, bronchial tree. B. Bronchopulmonary segments. Each bronchopulmonary segment is shaped like an irregular cone, with the apex at the origin of the segmental bronchus and the base projected peripherally onto the surface of the lung. A bronchopulmonary segment is the smallest functionally independent region of a lung and the smallest area of lung that can be isolated and removed without affecting adjacent regions. There are 10 bronchopulmonary segments in each lung, figure 3.48. Some of them fuse in the left lung. Pulmonary arteries. The right and left pulmonary arteries originate from the pulmonary trunk and carry deoxygenated blood to the lungs from the right ventricle of the heart, figure 3.49. The bifurcation of the pulmonary trunk occurs to the left of the midline, just inferior to vertebral level, TIV, and antero-inferiorly to the left of the bifurcation of the trachea, figure 3.4. 8 bronchopulmonary segments. A. Right lung. B. Left lung. Bronchopulmonary segments are numbered and named. 176. Right pulmonary artery. The right pulmonary artery is longer than the left and passes horizontally across the mediastinum, figure 3.49. It passes anteriorly and slightly inferiorly to the tracheal bifurcation and anteriorly to the right main bronchus and posteriorly to the ascending aorta, superior vena cava, and upper right pulmonary vein. The right pulmonary artery enters the root of the lung and gives off a large branch to the superior lobe of the lung. The main vessel continues through the hilum of the lung, gives off a second recurrent branch to the superior lobe, and then divides to supply the middle and inferior lobes. Left pulmonary artery. The left pulmonary artery is shorter than the right and lies anterior to the descending aorta and posterior to the superior pulmonary vein, figure 3.49. It passes through the root and hilum and branches within the lung. Pulmonary veins. On each side, a superior pulmonary vein and an inferior pulmonary vein carry oxygenated blood from the lungs back to the heart, figure 3.49. The veins begin at the hilum of the lung, pass through the root of the lung, and immediately drain into the left atrium. Bronchial arteries and veins. The bronchial arteries, figure 3.49, and veins constitute the nutritive vascular system of the pulmonary tissues. Bronchial walls and glands, walls of large vessels, and visceral pleura. They interconnect within the lung with branches of the pulmonary arteries and veins. The bronchial arteries originate from the thoracic aorta or one of its branches. A single right bronchial artery normally arises from the third posterior intercostal artery, but occasionally it originates from the upper left bronchial artery. 2 left bronchial arteries arise directly from the anterior surface of the thoracic aorta. The superior left bronchial artery arises at vertebral level TV, and the inferior one inferior to the left bronchus. The bronchial arteries run on the posterior surfaces of the bronchi and ramify in the lungs to supply pulmonary tissues. The bronchial veins drain into either the pulmonary veins or the left atrium and into the azygos vein on the right or into the superior intercostal vein or hemiazygos vein on the left. 3.49 pulmonary vessels. A. Diagram of an anterior view. B. Axial computed tomography image showing the left pulmonary artery branching from the pulmonary trunk. C. Axial computed tomography image just inferior to the image in B, showing the right pulmonary artery branching from the pulmonary trunk Innervation structures of the lung and the visceral pleura are supplied by visceral afferents and efferents distributed through the anterior pulmonary plexus and posterior pulmonary plexus, figure 3.50. These interconnected plexuses lie anteriorly and posteriorly to the tracheal bifurcation and main bronchi. The anterior plexus is much smaller than the posterior plexus. Branches of these plexuses, which ultimately originate from the sympathetic trunks and vagus nerves, are distributed along branches of the airway and vessels. Visceral efferents from monovagus nerves constrict the bronchioles. The sympathetic system dilates the bronchioles. Lymphatic drainage, superficial or subpleural, and deep lymphatics of the lung drain into lymph nodes called tracheobronchial nodes around the roots of lobar and main bronchi and along the sides of the trachea, figure 3.51. As a group, these lymph nodes extend from within the lung through the hilum and root and into the posterior mediastinum. Figure 3.50, pulmonary innervation. Figure 3.5, 1 lymphatic drainage of lungs. Efferent vessels from these nodes pass superiorly along the trachea to unite with similar vessels from parasternal nodes and brachiocephalic nodes, which are anterior to brachiocephalic veins in the superior mediastinum, to form the right and left bronchomediastinal trunks. These trunks drain directly into deep veins at the base of the neck, or may drain into the right lymphatic trunk or thoracic duct in the clinic. High-resolution lung CT, high-resolution computed tomography, HRCT, is a diagnostic method for assessing the lungs, but more specifically the interstitium of the lungs. The technique involves obtaining narrow cross-sectional slices of 1 to 2 millimeters. These scans enable the physician and radiologist to view the patterns of disease and their distribution. Diseases that may be easily demonstrated using this procedure include emphysema, figure 3.52, pneumoconiosis, coal workers' pneumoconiosis, and asbestosis. HRCT is also useful in regular follow-ups of patients with interstitial disease to monitor disease progression. In the clinic, imaging the lungs. Medical imaging of the lungs is important because they are one of the commonest sites for disease in the body. While the body is at rest, the lungs exchange up to 5 L of air per minute, and this may contain pathogens and other potentially harmful elements, e.g. allergens. Techniques to visualize the lung range from plain chest radiographs to high-resolution computed tomography, CT, which enables precise localization of a lesion within the lung in the clinic. Bronchoscopy. Patients who have an endobronchial lesion, i.e., a lesion within a bronchus, may undergo bronchoscopic evaluation of the trachea and its main branches, figure 3.53. The bronchoscope is passed through the nose into the oropharynx and is then directed by a control system past the vocal cords into the trachea. The bronchi are inspected and, if necessary, small biopsies are obtained. Bronchoscopy can also be used in combination with ultrasound, a technique known as EBUS, endobronchial ultrasound. An ultrasound probe is inserted through a working channel of the bronchoscope to visualize the airway walls and adjacent structures. EBUS allows an accurate localization of the lesion and therefore provides a higher diagnostic yield. It can be used for sampling of mediastinal and hilar lymph nodes or to assist in transbronchial biopsy of pulmonary nodules. Right main bronchus, figure 3.53, bronchoscopic evaluation. A, of the lower end of the trachea and its main branches. B, of tracheal bifurcation showing a tumor at the carina in the clinic. Lung cancer. It is important to stage lung cancer because the treatment depends on its stage. If a small malignant nodule is found within the lung, it can sometimes be excised and the prognosis is excellent. Unfortunately, many patients present with a tumor mass that has invaded structures in the mediastinum or the pleurae or has metastasized. The tumor may then be inoperable and is treated with radiotherapy and chemotherapy. Spread of the tumor is by lymphatics to lymph nodes within the ila, mediastinum, and root of the neck. A key factor affecting the prognosis and ability to cure the disease is the distant spread of metastases. Imaging methods to assess spread include plain radiography, figure 3.54a, computed tomography CT, figure 3.54bc, and magnetic resonance imaging MRI. Increasingly, radionuclide studies using fluorodeoxyglucose positron emission tomography, FDG-PET, figure 3.54d are being used. In FDG-PET, a gamma radiation emitter is attached to a glucose molecule. In areas of high metabolic activity, i.e. the tumor, excessive uptake occurs and is recorded by a gamma camera. Figure 3.54 imaging of the lungs. A. Standard posterior-anterior view of the chest showing tumor in upper right lung. B. Axial CT image of lungs showing tumor in right lung. C. Coronal CT image of lungs showing tumor in left lung extending into mediastinum. D. Radionuclide study using FDG-PET showing a tumor in the right lung. Mediastinum. The mediastinum is a broad central partition that separates the two laterally placed pleural cavities. Figure 3.55. It extends from the sternum to the bodies of the vertebrae and when from the superior thoracic aperture to the diaphragm. Figure 3.566. The mediastinum contains the thymus gland, the pericardial sac, the heart, the trachea, and the major arteries and veins. Additionally, the mediastinum serves as a passageway for structures such as the esophagus, thoracic duct, and various components of the nervous system as they traverse the thorax on their way to the abdomen. For organizational purposes, the mediastinum is subdivided into several smaller regions. A transverse plane extending from the sternal angle, the junction between the manubrium and the body of the sternum, to the intervertebral disc between vertebrae tib and TV separates the mediastinum into the superior mediastinum and inferior mediastinum, which is further partitioned into the anterior, middle, and posterior mediastinum by the pericardial sac. Figure 3.55 cross-section of the thorax showing the position of the mediastinum. The area anterior to the pericardial sac and posterior to the body of the sternum is the anterior mediastinum. The region posterior to the pericardial sac and the diaphragm and anterior to the bodies of the vertebrae is the posterior mediastinum. The area in the middle, which includes the pericardial sac and its contents, is the middle mediastinum, figure 3.57, anterior mediastinum. The anterior mediastinum is posterior to the body of the sternum and anterior to the pericardial sac. Figure 3.57. Its superior boundary is a transverse plane passing from the sternal angle to the intervertebral disc between vertebra tiv and TV, separating it from the superior mediastinum. Figure 3.57 subdivisions of the mediastinum. Its inferior boundary is the diaphragm. Laterally, it is bordered by the mediastinal part of parietal pleura on either side. The major structure in the anterior mediastinum is an inferior extension of the thymus gland, figure 3.58. Also present are fat, connective tissue, lymph nodes, mediastinal branches of the internal thoracic vessels, and sternopericardial ligaments, which pass from the posterior surface of the body of the sternum to the fibrous pericardium, middle mediastinum. The middle mediastinum is centrally located in the thoracic cavity. It contains the pericardium, heart, origins of the great vessels, various nerves, and smaller vessels. Pericardium. The pericardium is a fibroserous sac surrounding the heart and the roots of the great vessels. It consists of two components, the fibrous pericardium and the serous pericardium, figure 3.59. The fibrous pericardium is a tough connective tissue outer layer that defines the boundaries of the middle mediastinum. The serous pericardium is thin and consists of two parts. When parietal layer of serous pericardium lines the inner surface of the fibrous pericardium, the visceral layer epicardium of serous pericardium adheres to the heart and forms its outer covering. The parietal and visceral layers of serous pericardium are continuous at the roots of the great vessels. The narrow space created between the two layers of serous pericardium, containing a small amount of fluid, is the pericardial cavity. This potential space allows for the relatively uninhibited movement of the heart. Fibrous pericardium. The fibrous pericardium is a cone-shaped bag with its base on the diaphragm and its apex continuous with the adventitia, great vessels. Figure 3.59. The base is attached to the central tendon of the diaphragm into a small muscular area of the diaphragm on the left side. Anteriorly, it is attached to the posterior surface of the sternum by sternopericardial ligaments. These attachments help to retain the heart in its position in the thoracic cavity. The sake also limits cardiac distension. Figure 3.58 thymus. The phrenic nerves, which innervate the diaphragm and originate from spinal cord levels C3 to C5, pass through the fibrous pericardium and innervate the fibrous pericardium as they travel from their point of origin to their final destination. Figure 3.60. Their location within the fibrous pericardium is directly related to the embryological origin of the diaphragm and the changes that occur during the formation of the pericardial cavity. Similarly, the pericardiac phrenic vessels are also located within and supply the fibrous pericardium as they pass through the thoracic cavity. Serous pericardium. The parietal layer of serous pericardium is continuous with the visceral layer of serous pericardium around the roots of the great vessels. These reflections of serous pericardium, figure 3.61, occur in two locations, one superiorly surrounding the arteries, the aorta and the pulmonary trunk, a second more posteriorly surrounding the veins, the superior and inferior vena cava and the pulmonary veins. The zone of reflection surrounding the veins is J-shaped, and the cul-de-sac formed within the J, posterior to the left atrium, is the oblique pericardial sinus. A passage between the two sites of reflected serous pericardium is the transverse pericardial sinus. This sinus lies posterior to the ascending aorta and the pulmonary trunk, anterior to the superior vena cava, and superior to the left atrium. When the pericardium is opened anteriorly during surgery, a finger placed in the transverse sinus separates arteries from veins. A hand placed under the apex of the heart and moves superiorly slips into the oblique sinus, vessels, and nerves. The pericardium is supplied by branches from the internal thoracic, pericardiacophrenic, musculophrenic, and inferior phrenic arteries, and the thoracic aorta. Veins from the pericardium enter the azygos system of veins and the internal thoracic and superior phrenic veins. Nerves supplying the pericardium arise from the vagus nerve X, the sympathetic trunks, and the phrenic nerves. It is important to note that the source of somatic sensation, pain, from the parietal pericardium is carried by somatic afferent fibers in the phrenic nerves. For this reason, pain related to a pericardial problem may be referred to the supraclavicular region of the shoulder or lateral neck area dermatomes for spinal cord segments C3, C4, and C5, 188 figure. 3.6, one posterior portion of pericardial sac showing reflections of serous pericardium. In the clinic, pericarditis. Pericarditis is an inflammatory condition of the pericardium. Common causes are viral and bacterial infections, systemic illnesses, e.g., chronic renal failure, and after myocardial infarction. Pericarditis must be distinguished from myocardial infarction because the treatment and prognosis are quite different, as in patients with myocardial infarction. Patients in the clinic, pericardial effusion. Normally, only a tiny amount of fluid is present between the visceral and parietal layers of the serous pericardium. In certain situations, this space can be filled with excess fluid pericardial effusion, figure 3.62, because the fibrous pericardium is a relatively fixed structure that cannot expand easily. A rapid accumulation of excess fluid within the pericardial sac compresses the heart, cardiac tamponade, resulting in biventricular failure. Removing the fluid with a needle inserted into the pericardial sac can relieve the symptoms. With pericarditis, complain of continuous central chest pain that may radiate to one or both arms. Unlike myocardial infarction, however, the pain from pericarditis may be relieved by sitting forward. An electrocardiogram ECG is used to help differentiate between the two conditions. It usually shows diffuse ST elevation. Echocardiography can also be performed if there is clinical or radiographic suspicion of pericardial effusion. In the clinic, constrictive pericarditis, abnormal thickening of the pericardial sac, constrictive pericarditis, which usually involves only the parietal pericardium but can also less frequently involve the visceral layer, can compress the heart, impairing heart function, resulting in heart failure. It can present acutely but often results in a chronic condition when thickened pericardium with fibrin deposits causes pericardial inflammation, leading to chronic scarring and pericardial calcification. As a result, normal filling during the diastolic phase of the cardiac cycle is severely restricted. The diagnosis is made by inspecting the jugular venous pulse on the neck. In normal individuals, the jugular venous pulse drops on inspiration. In patients with constrictive pericarditis, the reverse happens, and this is called Kussmaul's sign. Treatment often involves surgical opening of the pericardial sac, heart, cardiac orientation. The general shape and orientation of the heart are that of a pyramid that has fallen over and is resting on one of its sides. Placed in the thoracic cavity, the apex of this pyramid projects forward, downward, and to the left, whereas the base is opposite the apex and faces in a posterior direction, figure 3.63. The sides of the pyramid consist of a diaphragmatic inferior surface on which the pyramid rests, an anterior sternocostal surface oriented anteriorly, and a right pulmonary surface and a left pulmonary surface, base, posterior surface, and apex. The base of the heart is quadrilateral and directed posteriorly. It consists of the left atrium, a small portion of the right atrium, and the proximal parts of the great veins, superior and inferior vena cavae, and the pulmonary veins, figure 3.64. Figure 3.6. 3 schematic illustration of the heart showing orientation, surfaces, and margins. Because the great veins enter the base of the heart, with the pulmonary veins entering the right and left sides of the left atrium, and the superior and inferior venae cavae at the upper and lower ends of the right atrium. The base of the heart is fixed posteriorly to the pericardial wall, opposite the bodies of vertebrae TV to TVI, TV to tics when standing. The esophagus lies immediately posterior to the base. From the base, the heart projects forward, downward, and to the left, ending in the apex. The apex of the heart is formed by the inferolateral part of the left ventricle, figure 3.65, and is positioned deep to the left fifth intercostal space, 8 to 9 centimeters from the midsternal line. Surfaces of the heart. The anterior surface faces anteriorly and consists mostly of the right ventricle, with some of the right atrium on the right and some of the left ventricle on the left, figure 3.65. The heart in the anatomical position rests on the diaphragmatic surface, which consists of the left ventricle and a small portion of the right ventricle, separated by the posterior interventricular groove, figure 3.66. This surface faces inferiorly, rests on the diaphragm, is separated from the base of the heart by the coronary sinus, and extends from the base to the apex of the heart. The left pulmonary surface faces the left lung, is broad and convex, and consists of the left ventricle and a portion of the left atrium, figure 3.66. The right pulmonary surface faces the right lung, is broad and convex, and consists of the right atrium, figure 3.66. Margins and borders. Some general descriptions of cardiac orientation refer to right, left, inferior, acute, and obtuse margins. And the right and left margins are the same as the right and left pulmonary surfaces of the heart. The inferior margin is defined as the sharp edge between the anterior and diaphragmatic surfaces of the heart, figs 3.63 and 3.65. It is formed mostly by the right ventricle and a small portion of the left ventricle near the apex. The obtuse margin separates the anterior and left pulmonary surfaces. Figure 3.63. It is round and extends from the left auricle to the cardiac apex. Figure 3.65. And is formed mostly by the left ventricle and superiorly by a small portion of the left auricle. For radiological evaluations, a thorough understanding of the structures defining the cardiac borders is critical. The right border in a standard posterior-anterior view consists of the superior vena cava, the right atrium, and the inferior vena cava, figure 3.67a. The left border in a similar view consists of the arch of the aorta, the pulmonary trunk, left auricle, and the left ventricle. The inferior border in this radiological study consists of the right ventricle and the left ventricle at the apex. In lateral views, the right ventricle is seen anteriorly, and the left atrium is visualized posteriorly, figure 3.67b. External sulci. Internal partitions divide the heart into 4 chambers, i.e. 2 atria and 2 ventricles, and produce surface or external grooves referred to as sulci. The coronary sulcus circles the heart, separating the atria from the ventricles, figure 3.68. As it circles the heart, it contains the right coronary artery, the small cardiac vein, the coronary sinus, and the circumflex branch of the left coronary artery. The anterior and posterior interventricular sulci separate the 2 ventricles. The anterior interventricular sulcus is on the anterior surface of the heart and contains the anterior interventricular artery and the great cardiac vein, and the posterior interventricular sulcus is on the diaphragmatic surface of the heart and contains the posterior interventricular artery and the middle cardiac vein. Figure 3.67 chest radiographs. A standard posterior-anterior view of the chest. B standard lateral view of the heart. These sulci are continuous inferiorly just to the right of the apex of the heart. Cardiac chambers. The heart functionally consists of 2 pumps separated by a partition, figure 3.69a. The right pump receives deoxygenated blood from the body and sends it to the lungs. The left pump receives oxygenated blood from the lungs and sends it to the body. Each pump consists of an atrium and a ventricle separated by a valve. The thin-walled atria receive blood coming into the heart, whereas the relatively thick-walled ventricles pump blood out of the heart. More force is required to pump blood through the body than through the lungs, so the muscular wall of the left ventricle is thicker than the right. Interatrial, interventricular, and atrioventricular septa separate the 4 chambers of the heart, figure 3.69b. The internal anatomy of each chamber is critical to its function. Figure 3.69a, the heart has 2 pumps. B, magnetic resonance image of mid-thorax showing all 4 chambers and septa, right atrium. In the anatomical position, the right border of the heart is formed by the right atrium. This chamber also contributes to the right portion of the heart's anterior surface. Blood returning to the right atrium enters through one of 3 vessels. These are the superior and inferior vena cavae, which together deliver blood to the heart from the body, and the coronary sinus, which returns blood from the walls of the heart itself. The superior vena cava enters the upper posterior portion of the right atrium, and the inferior vena cava and coronary sinus enter the lower posterior portion of the right atrium. From the right atrium, blood passes into the right ventricle through the right atrioventricular orifice. This opening faces forward and medially and is closed during ventricular contraction by the tricuspid valve. The interior of the right atrium is divided into 2 continuous spaces. Externally, this separation is indicated by a shallow vertical groove, the sulcus terminalis cordis, which extends from the right side of the opening of the superior vena cava to the right side of the opening of the inferior vena cava. Internally, this division is indicated by the crista terminalis, figure 3.70, which is a smooth muscular ridge that begins on the roof. of the atrium, just in front of the opening of the superior vena cava, and extends down the lateral wall to the anterior lip of the inferior vena cava. The space posterior to the crista is the sinus of vena cavae and is derived embryologically from the right horn of the sinus venosus. This component of the right atrium has smooth, thin walls, and both vena cavae empty into the space. The space anterior to the crista, including the right auricle, is sometimes referred to as the atrium proper. This terminology is based on its origin from the embryonic primitive atrium. Its walls are covered by ridges called the musculi pectinati, pectinate muscles, which fan out from the crista like the teeth of a comb. These ridges are also found in the right auricle, which is an ear-like, conical muscular pouch that externally overlaps the ascending aorta. An additional structure in the right atrium is the opening of the coronary sinus, which receives blood from most of the cardiac veins and opens medially to the opening of the inferior vena cava. Associated with these openings are small folds of tissue derived from the valve of the embryonic sinus venosus, the valve of the coronary sinus, and the valve of inferior vena cava, respectively. During development, the valve of the inferior vena cava helps direct incoming oxygenated blood through the foramen ovale and into the left atrium. Separating the right atrium from the left atrium is the interatrial septum, which faces forward and to the right because the left atrium lies posteriorly and to the left of the right atrium. A depression is clearly visible in the septum just above the orifice of the inferior vena cava. This is the fossa ovalis, oval fossa, with its prominent margin, the limbus fossa ovalis, border of the oval fossa. The fossa ovalis marks the location of the embryonic foramen ovale, which is an important part of fetal circulation. The foramen ovale allows oxygenated blood entering the right atrium through the inferior vena cava to pass directly to the left atrium and so bypass the lungs, which are non-functional before birth. Finally, numerous small openings, the openings of the smallest cardiac veins, the foramina of the venae cordis minime, are scattered along the walls of the right atrium. These are small veins that drain the myocardium directly into the right atrium. Right ventricle. In the anatomical position, the right ventricle forms most of the anterior surface of the heart and a portion of the diaphragmatic surface. The right atrium is to the right of the right ventricle, and the right ventricle is located in front of and to the left of the right atrioventricular orifice. Blood entering the right ventricle from the right atrium therefore moves in a horizontal and forward direction. The outflow tract of the right ventricle, which leads to the pulmonary trunk, is the conus arteriosus infundibulum. This area has smooth walls and derives from the embryonic bulbus cordis. The walls of the inflow portion of the right ventricle have numerous muscular irregular structures called trabeculae carneae, figure 3.71. Most of these are either attached to the ventricular walls throughout their length, forming ridges, or attached at both ends, forming bridges. A few trabeculae carneae papillary muscles have only one end attached to the ventricular surface, while the other end serves as the point of attachment for tendon-like fibrous cords, the chordae tendinae, which connect to the free edges of the cusps of the tricuspid valve. There are 3 papillary muscles in the right ventricle, named relative to their point of origin on the ventricular surface. They are the anterior, posterior, and septal papillary muscles. The anterior papillary muscle is the largest and most constant papillary muscle and arises from the anterior wall of the ventricle. The posterior papillary muscle may consist of 1, 2, or 3 structures, with some chordae tendinae arising directly from the ventricular wall. The septal papillary muscle is the most inconsistent papillary muscle, being either small or absent, with chordae tendinae emerging directly from the septal wall. A single specialized trabeculum, the septomarginal trabecula moderator band, forms a bridge between the lower portion of the interventricular septum and the base of the anterior papillary muscle. The septomarginal trabecula carries a portion of the cardiac conduction system, the right bundle of the atrioventricular bundle, to the anterior wall of the right ventricle. Tricuspid valve. The right atrioventricular orifice is closed during ventricular contraction by the tricuspid valve, right atrioventricular valve, so named because it usually consists of 3 cusps or leaflets. Figure 3.71. The base of each cusp is secured to the fibrous ring that surrounds the atrioventricular orifice. This fibrous ring helps to maintain the shape of the opening. The cusps are continuous with each other near their bases at sites termed commissures. The naming of the 3 cusps, the anterior, septal, and posterior cusps, is based on their relative position in the right ventricle. The free margins of the cusps are attached to the chordae tendineae, which arise from the tips of the papillary muscles. During filling of the right ventricle, the tricuspid valve is open, and the 3 cusps project into the right ventricle. Without the presence of a compensating mechanism, when the ventricular musculature contracts, the valve cusps would be forced upward with the flow of blood, and blood would move back into the right atrium. However, contraction of the papillary muscles attached to the cusps by chordae tendineae prevents the cusps from being everted into the right atrium. Simply put, the papillary muscles and associated chordae tendineae keep the valves closed during the dramatic changes in ventricular size that occur during contraction. In addition, chordae tendineae from 2 papillary muscles attached to each cusp. This helps prevent separation of the cusps during ventricular contraction. Proper closing of the tricuspid valve causes blood to exit the right ventricle and move into the pulmonary trunk. Necrosis of a papillary muscle following a myocardial infarction heart attack may result in prolapse of the related valve, is closed by the pulmonary valve, figure 371, which consists of 3 semilunar cusps, with free edges projecting upward into the lumen of the pulmonary trunk. The free superior edge of each cusp has a middle thickened portion, the nodule of the semilunar cusp, and a thin lateral portion, the lunula of the semilunar cusp, figure 3.72. At the apex of the infundibulum, the outflow tract of the right ventricle, the opening into the pulmonary trunk, pulmonary valve, the cusps are named the left, right, and anterior semilunar cusps. Relative to their fetal position before rotation of the outflow tracts from the ventricles is complete. Each cusp forms a pocket-like sinus, figure 372, a dilation in the wall of the initial portion of the pulmonary trunk. After ventricular contraction, the recoil of blood fills these pulmonary sinuses and forces the cusps closed. This prevents blood in the pulmonary trunk from refilling the right ventricle. Left atrium. The left atrium forms most of the base or posterior surface of the heart, figure 3.7. 2 posterior view of the pulmonary valve. As with the right atrium, the left atrium is derived embryologically from 2 structures. The posterior half or inflow portion receives the 4 pulmonary veins, figure 3.73. It has smooth walls and derives from the proximal parts of the pulmonary veins that are incorporated into the left atrium during development. And the anterior half is continuous with the left auricle. It contains musculi pectinati and derives from the embryonic primitive atrium. Unlike the crista terminalis in the right atrium, no distinct structure separates the 2 components of the left atrium. The interatrial septum is part of the anterior wall of the left atrium. The thin area or depression in the septum is the valve of the foramen ovale and is opposite the floor of the fossa ovalis in the right atrium. During development, the valve of the foramen ovale prevents blood from passing from the left atrium to the right atrium. This valve may not be completely fused in some adults, leaving a probe patent passage between the right atrium and the left atrium, left ventricle. The left ventricle lies anterior to the left atrium. It contributes to the anterior, diaphragmatic, and left pulmonary surfaces of the heart and forms the apex. Blood enters the ventricle through the left atrioventricular orifice and flows in a forward direction to the apex. The chamber itself is conical, is longer than the right ventricle, and has the thickest layer of myocardium. The outflow tract, the aortic vestibule, is posterior to the infundibulum of the right ventricle, has smooth walls, and is derived from the embryonic bulbous cordis. The trabeculi carneae in the left ventricle are fine and delicate in contrast to those in the right ventricle. The general appearance of the trabeculae with muscular ridges and bridges is similar to that of the right ventricle, figure 3.74. Papillary muscles, together with chordae tendini, are also observed, and their structure is as described above for the right ventricle. Two papillary muscles, the anterior and posterior papillary muscles, are usually found in the left ventricle and are larger than those of the right ventricle. In the anatomical position, the left ventricle is somewhat posterior to the right ventricle. The interventricular septum therefore forms the anterior wall and some of the wall on the right side of the left ventricle. The septum is described as having two parts, a muscular part and a membranous part. The muscular part is thick and forms the major part of the septum, whereas the membranous part is the thin upper part of the septum. A third part of the septum may be considered an atrioventricular part because of its position above the septal cusp of the tricuspid valve. This superior location places this part of the septum between the left ventricle and right atrium. Mitral valve. The left atrioventricular orifice opens into the posterior right side of the superior part of the left ventricle. It is closed during ventricular contraction by the mitral valve, left atrioventricular valve, which is also referred to as the bicuspid valve because it has two cusps, the anterior and posterior cusps, figure 3.74. The bases of the cusps are secured to a fibrous ring surrounding the opening, and the cusps are continuous with each other at the commissures. The coordinated action of the papillary muscles and chordae tendini is, as described for the right ventricle, figure 3.7. For internal view of the left ventricle, aortic valve. The aortic vestibule, or outflow tract of the left ventricle, is continuous superiorly with the ascending aorta. The opening from the left ventricle into the aorta is closed by the aortic valve. This valve is similar in structure to the pulmonary valve. It consists of three semilunar cusps, with the free edge of each projecting upward into the lumen of the ascending aorta, figure 3.5. Between the semilunar cusps and the wall of the ascending aorta are pocket-like sinuses, the right, left, and posterior aortic sinuses. The right and left coronary arteries originate from the right and left aortic sinuses. Because of this, the posterior aortic sinus and cusp are sometimes referred to as the non-coronary sinus and cusp. The functioning of the aortic valve is similar to that of the pulmonary valve with one important additional process. As blood recoils after ventricular contraction and fills the aortic sinuses, it is automatically forced into the coronary arteries because these vessels originate from the right and left aortic sinuses. Figure 3.75 anterior view of the aortic valve. In the clinic, valve disease. Valve problems consist of two basic types: incompetence insufficiency, which results from poorly functioning valves, and stenosis, a narrowing of the orifice caused by the valve's inability to open fully. Mitral valve disease is usually a mixed pattern of stenosis and incompetence, one of which usually predominates. Both stenosis and incompetence lead to a poorly functioning valve and subsequent heart changes, which include disappreciacular hypertrophy. This is appreciably less marked in patients with mitral stenosis, increased pulmonary venous pressure, and pulmonary edema, enlargement, dilation, and hypertrophy of the left atrium. Mitral valve stenosis can be congenital or acquired. In the latter, the most common cause is rheumatic fever. Stenosis usually occurs decades after an acute episode of rheumatic endocarditis. Aortic valve disease, both aortic stenosis and aortic regurgitation backflow, can produce marked heart failure. Aortic valve stenosis is the most common type of cardiac valve disease and results from atherosclerosis causing calcification of the valve leaflets. It can also be caused by post-inflammatory or post-traumatic conditions. These may lead to aortic regurgitation, such as infective endocarditis, degenerative valve disease, rheumatic fever, or trauma. Valve disease in the right side of the heart, affecting the tricuspid or pulmonary valve, is most likely caused by infection, intravenous drug use, alcoholism, indwelling catheters, and extensive burns predisposed to infection of the valves, particularly the tricuspid valve. The resulting valve dysfunction produces abnormal pressure changes in the right atrium and right ventricle, and these can induce cardiac failure. Cardiac skeleton. The cardiac skeleton is a collection of dense, fibrous connective tissue in the form of four rings with interconnecting areas in a plane between the atria and the ventricles. The four rings of the cardiac skeleton surround the two atrioventricular orifices, the aortic orifice, and opening of the pulmonary trunks. They are the annulus fibrosus. The interconnecting areas include the right fibrous trigone, which is a thickened area of connective tissue between the aortic ring and right atrioventricular ring, and the left fibrous trigone, which is a thickened area of connective tissue between the aortic ring and the left atrioventricular ring, figure 3.76. The cardiac skeleton helps maintain the integrity of the openings it surrounds and provides points of attachment for the cusps. It also separates the atrial musculature from the ventricular musculature. The atrial myocardium originates from the upper border of the rings, whereas the ventricular myocardium originates from the lower border of the rings. The cardiac skeleton also serves as a dense connective tissue partition that electrically isolates the atria from the ventricles. The atrioventricular bundle, which passes through the annulus, is the single connection between these two groups of myocardium. Coronary vasculature. Two coronary arteries arise from the aortic sinuses in the initial portion of the ascending aorta and supply the muscle and other tissues of the heart. They circle the heart in the coronary sulcus with marginal and interventricular branches in the interventricular sulci converging toward the apex of the heart, figure 3.77. The returning venous blood passes through cardiac veins, most of which empty into the coronary sinus. This large venous structure is located in the coronary sulcus on the posterior surface of the heart between the left atrium and left ventricle. The coronary sinus empties into the right atrium between the opening of the inferior vena cava and the right atrioventricular orifice. Coronary arteries. Right coronary artery. The right coronary artery originates from the right aortic sinus of the ascending aorta. It passes interiorly and then descends vertically in the coronary sulcus between the right atrium and right ventricle, figure 3.78a. On reaching the inferior margin of the heart, it turns posteriorly and continues in the sulcus onto the diaphragmatic surface and base of the heart. During this course, several branches arise from the main stem of the vessel. An early atrial branch passes in the groove between the right auricle and ascending aorta and gives off the sinuatrial nodal branch, figure 3.78a, which passes posteriorly around the superior vena cava to supply the sinuatrial node. A right marginal branch is given off as the right coronary artery approaches the inferior acute margin of the heart, figure 3.78ab, and continues along this border toward the apex of the heart. As the right coronary artery continues on the base diaphragmatic surface of the heart, it supplies a small branch to the atrioventricular node before, giving off its final major branch. The posterior interventricular branch, figure 3.78a, which lies in the posterior interventricular sulcus. The right coronary artery supplies the right atrium and right ventricle, the sinuatrial and atrioventricular nodes, the interatrial septum, a portion of the left atrium, the posterior-inferior 1/3 of the interventricular septum, and a portion of the posterior part of the left ventricle. Left coronary artery. The left coronary artery originates from the left aortic sinus of the ascending aorta. It passes between the pulmonary trunk and the left auricle before entering the coronary sulcus. Emerging from behind the pulmonary trunk, the artery divides into its two terminal branches, the anterior interventricular and the circumflex figure 3.78a. To the anterior interventricular branch, left anterior descending artery, LAD, figure 378ac, continues around the left side of the pulmonary trunk and descends obliquely toward the apex of the heart in the anterior interventricular sulcus, figure 3.78ac. During its course, one or two large diagonal branches may arise and descend diagonally across the anterior surface of the left ventricle. The circumflex branch, figure 3.78ac, courses toward the left in the coronary sulcus and onto the base diaphragmatic surface of the heart, and usually ends before reaching the posterior interventricular sulcus. A large branch, the left marginal artery, figure 378ac, usually arises from it and continues across the rounded obtuse margin of the heart. The distribution pattern of the left coronary artery enables it to supply most of the left atrium and left ventricle and most of the interventricular septum, including the atrioventricular bundle and its branches. Variations in the distribution patterns of coronary arteries. Several major variations in the basic distribution patterns of the coronary arteries occur. The distribution pattern described above for both right and left coronary arteries is the most common and consists of a right dominant coronary artery. This means that the posterior interventricular branch arises from the right coronary artery. The right coronary artery therefore supplies a large portion of the posterior wall of the left ventricle, and the circumflex branch of the left coronary artery is relatively small. 3.7 Cardiac vasculature. A. Anterior view. B. Superior view. Atria removed. Figure 3.78a. Anterior view of coronary arterial system, right dominant coronary artery. B. Left anterior oblique view of right coronary artery. C. Right anterior oblique view of left coronary artery. In contrast, in hearts with a left dominant coronary artery, the posterior interventricular branch arises from an enlarged circumflex branch and supplies most of the posterior wall of the left ventricle, figure 3. Another point of variation relates to the arterial supply to the sinuatrial and atrioventricular nodes. In most cases, these two structures are supplied by the right coronary artery. However, vessels from the circumflex branch of the left coronary artery occasionally supply these structures. In the clinic, clinical terminology for coronary arteries in practice, physicians use alternative names for the coronary vessels. The short left coronary artery is referred to as the left main stem vessel. One of its primary branches, the anterior interventricular artery, is termed the left anterior descending artery, LAD. Similarly, the terminal branch of the right coronary artery, the posterior interventricular artery, is termed the posterior descending artery, PDA. In the clinic, heart attack. A heart attack occurs when the perfusion to the myocardium is insufficient to meet the metabolic needs of the tissue, leading to irreversible tissue damage. The most common cause is a total occlusion of a major coronary artery. Coronary artery disease, occlusion of a major coronary artery, usually due to atherosclerosis, leads to inadequate oxygenation of an area of myocardium and cell death, figure 3.80. The severity of the problem will be related to the size and location of the artery involved, whether or not the blockage is complete, and whether there are collateral vessels to provide perfusion to the territory from other vessels. Depending on the severity, patients can develop pain, angina, or a myocardial infarction, MI, percutaneous coronary intervention. This is a technique in which a long, fine tube, a catheter, is inserted into the femoral artery in the thigh and passed through the external and common iliac arteries and into the abdominal aorta. It continues to be moved upward through the thoracic aorta to the origins of the coronary arteries. The coronaries may also be approached via the radial or brachial arteries. A fine wire is then passed into the coronary artery and is used across the stenosis. A fine balloon is then passed over the wire and may be inflated at the level of the obstruction, thus widening it. This is termed angioplasty. More commonly, this is augmented by placement of a fine wire mesh, a stent inside the obstruction to hold it open. Other percutaneous interventions are suction extraction of a coronary thrombus and rotary ablation of a plaque. Coronary artery bypass grafts. If coronary artery disease is too extensive to be treated by percutaneous intervention, surgical coronary artery bypass grafting may be necessary. The great saphenous vein in the lower limb is harvested and used as a graft. It is divided into several pieces, each of which is used to bypass blocked sections of the coronary arteries. The internal thoracic and radial arteries can also be used. Figure 3.8a and b, axial maximum intensity projection MIP-CT image through the heart. A, normal anterior interventricular left anterior descending artery. B, stenotic calcified anterior interventricular left anterior descending artery. C and D, vertical long axis multiplanar reformation MRP-CT image through the heart. C, normal anterior interventricular left anterior descending artery. D, stenotic calcified anterior interventricular left anterior descending artery in the clinic. Classic symptoms of heart attack. The typical symptoms are chest heaviness or pressure, which can be severe, lasting more than 20 minutes and often associated with sweating. The pain in the chest, which may be described as an elephant sitting on my chest, or by using a clenched fist to describe. The pain Levine sign often radiates to the arms, left more common than the right, and can be associated with nausea. The severity of ischemia and infarction depends on the rate at which the occlusion or stenosis has occurred, and whether or not collateral channels have had a chance to develop. In the clinic, common congenital heart defects. The most common abnormalities that occur during development are those produced by a defect in the atrial and ventricular septa. A defect in the interatrial septum allows blood to pass from one side of the heart to the other from the chamber, with the higher pressure to the chamber. With the lower pressure, this is clinically referred to as a shunt. An atrial septal defect, ASD, allows oxygenated blood to flow from the left atrium, higher pressure across the ASD into the right atrium, lower pressure, resulting in a left to right shunt and volume overload in the right-sided circulation. Many patients with ASD are asymptomatic, but in some cases the ASD may cause symptoms and needs to be closed surgically or by endovascular devices. Occasionally, increased blood flow into the right atrium over many years leads to right atrial and right ventricular hypertrophy and enlargement of the pulmonary trunk, resulting in pulmonary arterial hypertension. In such cases, the patients can present with shortness of breath, increasing tiredness, palpitations, fainting episodes, and heart failure. In ASD, the left ventricle is not enlarged as it is not affected by increased returning blood volume. The most common of all congenital heart defects are those that occur in the ventricular septum. Ventriculoseptal defect, VSD. These lesions are most frequent in the membranous portion of the septum, and they allow blood to flow from the left ventricle, higher pressure to the right ventricle, lower pressure, leading to an abnormal communication between the systemic and pulmonary circulation. This leads to right ventricular hypertrophy, increased pulmonary blood flow, elevated arterial pulmonary pressure, and increased blood volume returning to the left ventricle, causing its dilation. Increased pulmonary pressure in most severe cases may cause pulmonary edema. If large enough and left untreated, VSDs can produce marked clinical problems that might require surgery. VSD may be an isolated abnormality or part of a syndromic constellation, such as the tetralogy of Fallot. In the clinic, are heart attack symptoms the same in men and women? Although men and women can experience the typical symptoms of severe chest pain, cold sweats, and pain in the left arm, women are more likely than men to have subtler, less recognizable symptoms. These may include abdominal pain, achiness in the jaw or back, nausea, shortness of breath, or simply fatigue. The mechanism of this difference is not understood, but it is important to consider cardiac ischemia for a wide range of symptoms. The tetralogy of Fallot, the most common cyanotic congenital heart disorder diagnosed soon after birth, classically consists of 4 abnormalities: pulmonary stenosis, VSD, overriding aorta, originating to a varying degree from the right ventricle, and right ventricular hypertrophy. The underdevelopment of the right ventricle and pulmonary stenosis reduce blood flow to the lungs, leading to reduced volume of oxygenated blood returning to the heart. The defect in the interventricular septum causes mixing of oxygenated and non-oxygenated blood. The mixed blood is then delivered by the aorta to the major organs, resulting in poor oxygenation and cyanosis. Infants can present with cyanosis at birth or develop episodes of cyanosis while feeding or crying, TET spells. Most affected infants require surgical intervention. The advent of cardiopulmonary bypass was crucial in delivering highly satisfactory surgical results. Occasionally, the ductus arteriosus, which connects the left branch of the pulmonary artery to the inferior aspect of the aortic arch, fails to close at birth. This is termed a patent or persistent ductus arteriosus, PDA. When this occurs, the oxygenated blood in the aortic arch, higher pressure, passes into the left branch of the pulmonary artery, lower pressure, and produces pulmonary hypertension and left atrial and ventricular enlargement. The prognosis in patients with isolated PDA is extremely good, as most do not have any major sequelae after surgical closure. All of these defects produce a left-to-right shunt, indicating that oxygenated blood from the left side of the heart is being mixed with deoxygenated blood from the right side of the heart before being recirculated into the pulmonary circulation. These shunts are normally compatible with life, but surgery or endovascular treatment may be necessary. Rarely a shunt is right to left. In isolation, this is fatal, however. This type of shunt is often associated with other anomalies, so some deoxygenated blood is returned to the lungs and the systemic circulation. In the clinic, cardiac auscultation. Auscultation of the heart reveals the normal audible cardiac cycle, which allows the clinician to assess heart rate, rhythm, and regularity. Furthermore, cardiac murmurs that have characteristic sounds within the phases of the cardiac cycle can be demonstrated. Figure 3.81. Figure 3.81. Heart sounds and how they relate to valve closure, the electrocardiogram, ECG, and ventricular pressure. Cardiac veins. The coronary sinus receives 4 major tributaries: the great, middle, small, and posterior cardiac veins. Great cardiac vein. The great cardiac vein begins at the apex of the heart, figure 3.82a. It ascends in the anterior interventricular sulcus, where it is related to the anterior interventricular artery and is often termed the anterior interventricular vein. Reaching the coronary sulcus, the great cardiac vein turns to the left and continues onto the base diaphragmatic surface of the heart. At this point, it is associated with the circumflex branch of the left coronary artery, continuing along its path in the coronary sulcus. The great cardiac vein gradually enlarges to form the coronary sinus, which enters the right atrium, figure 3.82b. Middle cardiac vein. The middle cardiac vein, posterior interventricular vein, begins near the apex of the heart and ascends in the posterior interventricular sulcus toward the coronary sinus, figure 3.82b. It is associated with the posterior interventricular branch of the right or left coronary artery throughout its course. Small cardiac vein. The small cardiac vein begins in the lower anterior section of the coronary sulcus between the right atrium and right ventricle, figure 3.82a. It continues in this groove onto the base diaphragmatic surface of the heart, where it enters the coronary sinus at its atrial end. It is a companion of the right coronary artery throughout its course and may receive the right marginal vein, figure 3.82a. This small vein accompanies the marginal branch of the right coronary artery along the acute margin of the heart. If the right marginal vein does not join the small cardiac vein, it enters the right atrium directly, posterior cardiac vein. The posterior cardiac vein lies on the posterior surface of the left ventricle just to the left of the middle cardiac vein, figure 3.82b. It either enters the coronary sinus directly or joins the great cardiac vein. Other cardiac veins. 2 additional groups of cardiac veins are also involved in the venous drainage of the heart. The anterior veins of the right ventricle, anterior cardiac veins, are small veins that arise on the anterior surface of the right ventricle. Figure 3.82a. They cross the coronary sulcus and enter the anterior wall of the right atrium. They drain the anterior portion of the right ventricle. The right marginal vein may be part of this group if it does not enter the small cardiac vein. A group of smallest cardiac veins, venae cordis minime, or veins of Thebesius, have also been described, draining directly into the cardiac chambers. They are numerous in the right atrium and right ventricle, are occasionally associated with the left atrium, and are rarely associated with the left ventricle. Coronary lymphatics. The lymphatic vessels of the heart follow the coronary arteries and drain mainly into unbrachiocephalic nodes anterior to the brachiocephalic veins and tracheobronchial nodes at the inferior end of the trachea. Figure 3.8. 2 major cardiac veins. A. Anterior view of major cardiac veins. B. Posterior inferior view of major cardiac veins. Cardiac conduction system. The musculature of the atria and ventricles is capable of contracting spontaneously. The cardiac conduction system initiates and coordinates contraction. The conduction system consists of nodes and networks of specialized cardiac muscle cells organized into 4 basic components: the sinuatrial node, the atrioventricular node, the atrioventricular bundle with its right and left bundle branches, and subendocardial plexus of conduction cells, the Purkinje fibers. The unique distribution pattern of the cardiac conduction system establishes an important unidirectional pathway of excitation-contraction. Throughout its course, large branches of the conduction system are insulated from the surrounding myocardium by connective tissue. This tends to decrease inappropriate stimulation and contraction of cardiac muscle fibers. The number of functional contacts between the conduction pathway and cardiac musculature greatly increases in the subendocardial network. Thus, a unidirectional wave of excitation and contraction is established, which moves from the papillary muscles and apex of the ventricles to the arterial outflow tracts. In the clinic, cardiac conduction system. The cardiac conduction system can be affected by coronary artery disease. The normal rhythm may be disturbed if the blood supply to the coronary conduction system is disrupted. If a dysrhythmia affects the heart rate or the order in which the chambers contract, heart failure and death may ensue. Sinuatrial node. Impulses begin at the sinuatrial node, the cardiac pacemaker. This collection of cells is located at the superior end of the crista terminalis, at the junction of the superior vena cava and the right atrium, figure 3.83a. This is also the junction between the parts of the right atrium derived from the embryonic sinus venosus and the atrium proper. The excitation signals generated by the sinuatrial node spread across the atria, causing the muscle to contract. Atrioventricular node. Concurrently, the wave of excitation in the atria stimulates the atrioventricular node, which is located near the opening of the coronary sinus, close to the attachment of the septal cusp of the tricuspid valve, and within the atrioventricular septum, figure 3.83a. The atrioventricular node is a collection of specialized cells that forms the beginning of an elaborate system of conducting tissue, the atrioventricular bundle, which extends the excitatory impulse to all ventricular musculature. Atrioventricular bundle. The atrioventricular bundle is a direct continuation of the atrioventricular node, figure 3.83a. It follows along the lower border of the membranous part of the interventricular septum before splitting into right and left bundles. The right bundle branch continues on the right side of the interventricular septum toward the apex of the right ventricle. From the septum, it enters the septomarginal trabecula to reach the base of the anterior papillary muscle. At this point, it divides and is continuous with the final component of the cardiac conduction system, the subendocardial plexus of ventricular conduction cells or Purkinje fibers. This network of specialized cells spreads throughout the ventricle to supply the ventricular musculature, including the papillary muscles. The left bundle branch passes to the left side of the muscular interventricular septum and descends to the apex of the left ventricle, figure 3.83b. Along its course, it gives off branches that eventually become continuous with the subendocardial plexus of conduction cells, Purkinje fibers. As with the right side, this network of specialized cells spreads the excitation impulses throughout the left ventricle. Cardiac innervation. The autonomic division of the peripheral nervous system is directly responsible for regulating in heart rate on force of each contraction and in cardiac output. Branches from both the parasympathetic and sympathetic systems contribute to the formation of the cardiac plexus. This plexus consists of a superficial part inferior to the aortic arch and between it and the pulmonary trunk, figure 3.84a, and a deep part between the aortic arch and the tracheal bifurcation, figure 3.84b. From the cardiac plexus, small branches that are mixed nerves containing both sympathetic and parasympathetic fibers supply the heart. These branches affect nodal tissue and other components of the conduction system, coronary blood vessels, and atrial and ventricular musculature, figure 3.8, for cardiac plexus. A, superficial. B, deep. Parasympathetic innervation. Stimulation of the parasympathetic system and increases heart rate, induces force of contraction, and constricts the coronary arteries. The preganglionic parasympathetic fibers reach the heart as cardiac branches from the right and left vagus nerves. They enter the cardiac plexus and synapse and ganglia, located either within the plexus or in the walls of the atria. Sympathetic innervation. Stimulation of the sympathetic system increases heart rate and increases the force of contraction. Sympathetic fibers reach the cardiac plexus through the cardiac nerves from the sympathetic trunk. Preganglionic sympathetic fibers from the upper 4 or 5 segments of the thoracic spinal cord enter and move through the sympathetic trunk. They synapse in cervical and upper thoracic sympathetic ganglia, and postganglionic fibers proceed as bilateral branches from the sympathetic trunk to the cardiac plexus. Visceral afferents. Visceral afferents from the heart are also a component of the cardiac plexus. These fibers pass through the cardiac plexus and return to the central nervous system in the cardiac nerves from the sympathetic trunk and in the vagal cardiac branches. The afferents associated with the vagal cardiac nerves return to the vagus nerve X. They sense alterations in blood pressure and blood chemistry and are therefore primarily concerned with cardiac reflexes. The afferents associated with the cardiac nerves from the sympathetic trunks return to either the cervical or the thoracic portions of the sympathetic trunk. If they are in the cervical portion of the trunk, they normally descend to the thoracic region, where they re-enter the upper 4 or 5 thoracic spinal cord segments, along with the afferents from the thoracic region of the sympathetic trunk. Visceral afferents associated with the sympathetic system conduct pain sensation from the heart, which is detected at the cellular level as tissue-damaging events, i.e. cardiac ischemia. This pain is often referred to cutaneous regions supplied by the same spinal cord levels. See in the clinic, referred pain, P46 in case 1, PP 244 to 246. Pulmonary trunk. The pulmonary trunk is contained within the pericardial sac. Figure 3.85 is covered by the visceral layer of cirrus. pericardium and is associated with the ascending aorta in a common sheath. It arises from the conus arteriosus of the right ventricle at the opening of the pulmonary trunk slightly anterior to the aortic orifice and ascends, moving posteriorly and to the left, lying initially anterior and then to the left of the ascending aorta at approximately the level of the intervertebral disc between vertebrae TV and TVI, opposite the left border of the sternum posterior to the third left costal cartilage. The pulmonary trunk divides into the right pulmonary artery, which passes to the right posterior to the ascending aorta, and the superior vena cava to enter the right lung, and the left pulmonary artery, which passes inferiorly to the arch of the aorta and anteriorly to the descending aorta to enter the left lung, ascending aorta. The ascending aorta is contained within the pericardial sac and is covered by a visceral layer of serous pericardium, which also surrounds the pulmonary trunk in a common sheath, figure 3.85a. The origin of the ascending aorta is the aortic orifice at the base of the left ventricle, which is level with the lower edge of the third left costal cartilage, posterior to the left half of the sternum, moving superiorly, slightly forward into the right. The ascending aorta continues to the level of the second right costal cartilage. At this point, it enters the superior mediastinum and is then referred to as the arch of the aorta. Immediately superior to the point where the ascending aorta arises from the left ventricle are three small outward bulges opposite the semilunar cusps of the aortic valve. These are the posterior right and left aortic sinuses. The right and left coronary arteries originate from the right and left aortic sinuses, respectively. Other vasculature. The inferior half of the superior vena cava is located within the pericardial sac, figure 3.85b. It passes through the fibrous pericardium at approximately the level of the second costal cartilage and enters the right atrium at the lower level of the third costal cartilage. The portion within the pericardial sac is covered with serous pericardium except for a small area on its posterior surface. After passing through the diaphragm at approximately the level of vertebra TVE, the inferior vena cava enters the fibrous pericardium. A short portion of this vessel is within the pericardial sac before entering the right atrium. While within the pericardial sac, it is covered by serous pericardium, except for a small portion of its posterior surface, figure 3.85b. A very short segment of each of the pulmonary veins is also within the pericardial sac. These veins, usually two from each lung, pass through the fibrous pericardium and enter the superior region of the left atrium on its posterior surface. In the pericardial sac, all but a portion of the posterior surface of these veins is covered by serous pericardium. In addition, the oblique pericardial sinus is between the right and left pulmonary veins. Within the pericardial sac, figure 3.85b. Superior mediastinum. The superior mediastinum is posterior to the manubrium of the sternum and anterior to the bodies of the first four thoracic vertebrae, see figure 3.57. Its superior boundary is an oblique plane passing from the jugular notch upward and posteriorly to the superior border of vertebra TI. Inferiorly, a transverse plane passing from the sternal angle to the intervertebral disc between vertebra tiv separates it from the inferior mediastinum. Laterally, it is bordered by the mediastinal part of the parietal pleura on either side. The superior mediastinum is continuous with the neck above and with the inferior mediastinum below. The major structures found in the superior mediastinum, figs 3, include thymus, right and left brachiocephalic veins, and left superior intercostal vein, superior vena cava, arch of the aorta with its three large branches, trachea, esophagus, phrenic nerves, and vagus nerves, in left recurrent laryngeal branch of the left vagus nerve, thoracic duct and other small nerves, blood vessels, and lymphatics. Thymus. The thymus is the most anterior component of the superior mediastinum, lying immediately posterior to the manubrium of the sternum. It is an asymmetrical bilobe structure, see figure 3.58. The upper extent of the thymus can reach into the neck as high as the thyroid gland. A lower portion typically extends into the anterior mediastinum over the pericardial sac. Involved in the early development of the immune system, the thymus is a large structure in the child, begins to atrophy after puberty, and shows considerable size variation in the adult. In the elderly adult, it is barely identifiable as an organ, consisting mostly of fatty tissue that is sometimes arranged as two lobulated fatty structures. Arteries to the thymus consist of small branches originating from the internal thoracic arteries. Venous drainage is usually into the left brachiocephalic vein and possibly into the internal thoracic veins. Lymphatic drainage returns to multiple groups of nodes at one or more of the following locations: along the internal thoracic arteries peristernal, metatracheal bifurcation, tracheobronchial, and in the root of the neck, in the clinic. Ectopic parathyroid glands in the thymus. The parathyroid glands develop from the third pharyngeal pouch, which also forms the thymus. The thymus is therefore a common site for ectopic parathyroid glands and, potentially, ectopic parathyroid hormone production. Right and left brachiocephalic veins. The left and right brachiocephalic veins are located immediately posterior to the thymus. They form on each side at the junction between the internal jugular and subclavian veins, see figure 3.86. The left brachiocephalic vein crosses the midline and joins with the right brachiocephalic vein to form the superior vena cava, figure 3.88. The right brachiocephalic vein begins posterior to the medial end of the right clavicle and passes vertically downward, forming the superior vena cava when it is joined by the left brachiocephalic vein. Venous tributaries include the vertebral, first posterior intercostal, and internal thoracic veins. The inferior thyroid and thymic veins may also drain into it. The left brachiocephalic vein begins posterior to the medial end of the left clavicle. It crosses to the right, moving in a slightly inferior direction, and joins with the right brachiocephalic vein to form the superior vena cava posterior to the lower edge of the right first costal cartilage close to the right sternal border. Venous tributaries include the vertebral, first posterior intercostal, left superior intercostal, inferior thyroid, and internal thoracic veins. It may also receive thymic and pericardial veins. The left brachiocephalic vein crosses the midline posterior to the manubrium in the adult. In infants and children, the left brachiocephalic vein rises above the superior border of the manubrium and therefore is less protected. Left superior intercostal vein. The left superior intercostal vein receives the second, third, and sometimes the fourth posterior intercostal veins, usually the left bronchial veins and sometimes the left pericardiophrenic vein. It passes over the left side of the aortic arch, lateral to the left vagus nerve and medial to the left phrenic nerve, before entering the left brachiocephalic vein, figure 3.89. Inferiorly, it may connect with the accessory hemiazygos vein, superior hemiazygos vein, figure 3.8, left superior intercostal vein, superior vena cava. The vertically oriented superior vena cava begins posterior to the lower edge of the right first costal cartilage, where the right and left brachiocephalic veins join, and terminates at the lower edge of the right third costal cartilage, where it joins the right atrium, see figure 3.86. The lower half of the superior vena cava is within the pericardial sac and is therefore contained in the middle mediastinum. The superior vena cava receives the azygos vein immediately before entering the pericardial sac and may also receive pericardial and mediastinal veins. The superior vena cava can be easily visualized, forming part of the right superlateral border of the mediastinum on a chest radiograph, see figure 3.67a. In the clinic, venous access for central and dialysis lines. Large systemic veins are used to establish central venous access for administering large amounts of fluid, drugs, and blood. Most of these lines, small bore tubes, are introduced through venous puncture into the axillary, subclavian, or internal jugular veins. The lines are then passed through the main veins of the superior mediastinum, with the tips of the lines usually residing in the distal portion of the superior vena cava or in the right atrium. Similar devices, such as dialysis lines, are inserted into patients who have renal failure so that a large volume of blood can be aspirated through one channel and reinfused through a second channel in the clinic, using the superior vena cava to access the inferior vena cava. Because the superior and inferior venae cavae are oriented along the same vertical axis, a guide wire, catheter, or line can be passed from the superior vena cava through the right atrium and into the inferior vena cava. This is a common route of access for such procedures as transjugular liver biopsy, transjugular intrahepatic portosystemic shunt tips, and insertion of an inferior vena cava filter to catch emboli dislodged from veins in the lower limb and pelvis, i.e. patients with deep vein thrombosis DVT, arch of aorta and its branches. The thoracic portion of the aorta can be divided into ascending aorta, arch of the aorta, and thoracic descending aorta. Only the arch of the aorta is in the superior mediastinum. It begins when the ascending aorta emerges from the pericardial sac and courses upward, backward, and to the left as it passes through the superior mediastinum, ending on the left side at vertebral level tiv. See figure 3.86, extending as high as the mid-level of the manubrium of the sternum. The arch is initially anterior and finally lateral to the trachea. 3 branches arise from the superior border of the arch of the aorta. At their origins, all 3 are crossed anteriorly by the left brachiocephalic vein. The first branch. Beginning on the right, the first branch of the arch of the aorta is the brachiocephalic trunk, figure 3.90. It is the largest of the 3 branches, and at its point of origin behind the manubrium of the sternum is slightly anterior to the other 2 branches. It ascends slightly posteriorly and to the right. At the level of the upper edge of the right sternoclavicular joint, the brachiocephalic trunk divides into the right common carotid artery and the right subclavian artery. See figure 3.86. The arteries mainly supply the right side of the head and neck and the right upper limb, respectively. Occasionally, the brachiocephalic trunk has a small branch, the thyroid ima artery, which contributes to the vascular supply of the thyroid gland. The second branch of the arch of the aorta, is the left common carotid artery, figure 3.90. It arises from the arch immediately to the left and slightly posterior to the brachiocephalic trunk and ascends through the superior mediastinum along the left side of the trachea. The left common carotid artery supplies the left side of the head and neck. The third branch of the arch of the aorta is the left subclavian artery, figure 3.90. It arises from the arch of the aorta immediately to the left of and slightly posterior to the left common carotid artery and ascends through the superior mediastinum along the left side of the trachea. The left subclavian artery is the major blood supply to the left upper limb. Ligamentum arteriosum. The ligamentum arteriosum is also in the superior mediastinum and is important in embryonic circulation when it is a patent vessel, the ductus arteriosus. It connects the pulmonary trunk with the arch of the aorta and allows blood to bypass the lungs during development, figure 3.90. The vessel closes soon after birth and forms the ligamentous connection observed in the adult, figure 3.90, superior mediastinum with thymus and venous channels removed. In the clinic, coarctation of the aorta. Coarctation of the aorta is a congenital abnormality in which the aortic lumen is constricted just distal to the origin of the left subclavian artery. At this point, the aorta becomes significantly narrowed, and the blood supply to the lower limbs and abdomen is diminished. Over time, collateral vessels develop around the chest wall and abdomen to supply the lower body. Dilated and tortuous intercostal. In the clinic, thoracic aorta, diffuse atherosclerosis of the thoracic aorta may occur in patients with vascular disease, but this rarely produces symptoms. There are, however, two clinical situations in which aortic pathology can produce life-threatening situations. Trauma. The aorta has three fixed points of attachment: the aortic valve, the ligamentum arteriosum, and the point of passing behind the median arcuate ligament of the diaphragm to enter the abdomen. The rest of the aorta is relatively free from attachment to other structures of the mediastinum. A serious deceleration injury, e.g., in a road traffic accident, is most likely to cause aortic trauma at these fixed points. Aortic dissection. In certain conditions, such as in severe arteriovascular disease, the wall of the aorta can split longitudinally, creating a false channel which may or may not rejoin into the true lumen distally, figure 3.91. This aortic dissection occurs between the intima and media anywhere along its length. If, in the clinic, aortic arch and its anomalies, the normal aortic arch courses to the left of the trachea and passes over the left main bronchus. A right-sided aortic arch occurs when the vessel courses to the right of the trachea and passes over the right main bronchus. A right-sided arch of aorta is rare and may be asymptomatic. It can be associated with dextrocardia right-sided heart, and in some instances with complete situs inversus left-to-right inversion of the body's organs. It can also be associated with abnormal branching of the great vessels, particularly with an aberrant left subclavian artery. Vessels, which form a bypass to supply the descending thoracic aorta, may lead to erosions of the inferior margins of the ribs. This can be appreciated on chest radiographs as inferior rib notching and is usually seen in long-standing cases. The coarctation also affects the heart, which has to pump the blood at higher pressure to maintain peripheral perfusion. This in turn may produce cardiac failure. It occurs in the ascending aorta or arch of the aorta. Blood flow in the coronary and cerebral arteries may be disrupted, resulting in myocardial infarction or stroke. In the abdomen, the visceral vessels may be disrupted, producing ischemia to the gut or kidneys. Figure 3.9, one axial CT showing aortic dissection in the clinic. Abnormal origin of great vessels. Great vessels occasionally have an abnormal origin, including and a common origin of the brachiocephalic trunk and the left common carotid artery, the left vertebral artery originating from the aortic arch, and the right subclavian artery originating from the distal portion of the aortic arch and passing behind the esophagus to supply the right arm. As a result, the great vessels form a vascular ring around the trachea and the esophagus, which can potentially produce difficulty swallowing. This configuration is one of the most common aortic arch abnormalities. Trachea and esophagus. The trachea is a midline structure that is palpable in the jugular notch as it enters the superior mediastinum. Posterior to it is the esophagus, which is immediately anterior to the vertebral column, figure 3.92 and see figs 3.86 and 3.87. Significant mobility exists in the vertical positioning of these structures as they pass through the superior mediastinum. Swallowing and breathing cause positional shifts, as may disease and the use of specialized instrumentation. As the trachea and esophagus pass through the superior mediastinum, they are crossed laterally by the azygos vein on the right side and the arch of the aorta on the left side. The trachea divides into the right and left main bronchi at, or just inferior to, the transverse plane between the sternal, angle and vertebral level TIV, figure 3.93, whereas the esophagus continues into the posterior mediastinum. Nerves of the superior mediastinum, vagus nerves. The vagus nerves X pass through the superior and posterior divisions of the mediastinum on their way to the abdominal cavity. As they pass through the thorax, they provide parasympathetic innervation to the thoracic viscera and carry visceral afferents from the thoracic viscera, thorax. Visceral afferents in the vagus nerves relay information to the central nervous system about normal physiological processes and reflex activities. They do not transmit pain sensation. Right vagus nerve. The right vagus nerve enters the superior mediastinum and lies between the right brachiocephalic vein and the brachiocephalic trunk. It descends in a posterior direction toward the trachea, figure 3.94, crosses the lateral surface of the trachea, and passes posteriorly to the root of the right lung to reach the esophagus. Just before the esophagus, it is crossed by the arch of the azygos vein. As the right vagus nerve passes through the superior mediastinum, it gives branches to the esophagus, cardiac plexus, and pulmonary plexus. Left vagus nerve. The left vagus nerve enters the superior mediastinum posterior to the left brachiocephalic vein and between the left common carotid and left subclavian arteries, figure 3.95. As it passes into the superior mediastinum, it lies just deep to the mediastinal part of the parietal pleura and crosses the left side of the arch of the aorta. It continues to descend in a posterior direction and passes posterior to the root of the left lung to reach the esophagus in the posterior mediastinum. As the left vagus nerve passes through the superior mediastinum, it gives branches to the esophagus, the cardiac plexus, and the pulmonary plexus. The left vagus nerve also gives rise to the left recurrent laryngeal nerve, which arises from it at the inferior margin of the arch of the aorta just lateral to the ligamentum arteriosum. The left recurrent laryngeal nerve passes inferior to the arch of the aorta before ascending on its medial surface. Entering a groove between the trachea and esophagus, the left recurrent laryngeal nerve continues superiorly to enter the neck and terminate in the larynx, figure 3.96, phrenic nerves. The phrenic nerves arise in the cervical region mainly from the fourth, but also from the third and fifth cervical spinal cord segments. The phrenic nerves descend through the thorax to supply motor and sensory innervation to the diaphragm and its associated membranes. As they pass through the thorax, they provide innervation through somatic afferent fibers to the mediastinal pleura, fibrous pericardium, and parietal layer of serous pericardium. Right phrenic nerve. The right phrenic nerve enters the superior mediastinum lateral to the right vagus nerve and lateral and slightly. Figure 3.96, left recurrent laryngeal nerve passing through the superior mediastinum posterior to the beginning of the right brachiocephalic vein. See figure 3.94. It continues inferiorly along the right side of this vein and the right side of the superior vena cava. On entering the middle mediastinum, the right phrenic nerve descends along the right side of the pericardial sac, within the fibrous pericardium, anterior to the root of the right lung. The pericardiophrenic vessels accompany it through most of its course. In the thorax, see figure 3.60. It leaves the thorax by passing through the diaphragm with the inferior vena cava. Left phrenic nerve. The left phrenic nerve enters the superior mediastinum in a position similar to the path taken by the right phrenic nerve. It lies lateral to the left vagus nerve and lateral and slightly posterior to the beginning of the left brachiocephalic vein. See figure 3.9, and continues to descend across the left lateral surface of the arch of the aorta, passing superficially to the left vagus nerve and the left superior intercostal vein. On entering the middle mediastinum, the left phrenic nerve follows the left side of the pericardial sac within the fibrous pericardium anterior to the root of the left lung and is accompanied by the pericardiophrenic vessels. See figure 3.60. It leaves the thorax by piercing the diaphragm near the apex of the heart. In the clinic, the vagus nerves, recurrent laryngeal nerves, and hoarseness, the left recurrent laryngeal nerve, is a branch of the left vagus nerve. It passes between the pulmonary artery and the aorta, a region known clinically as the aortopulmonary window, and may be compressed in any patient with a pathological mass in this region. This compression results in left vocal cord paralysis and hoarseness of the voice. Lymph node enlargement, often associated with the spread of lung cancer, is a common condition that may produce compression. Chest radiography is therefore usually carried out for all patients whose symptoms include a hoarse voice. More superiorly, in the root of the neck, the right vagus nerve gives off the right recurrent laryngeal nerve, which hooks around the right subclavian artery as it passes over the cervical pleura. If a patient has a hoarse voice and a right vocal cord palsy is demonstrated laryngoscopy, chest radiography with an apical lordotic view should be obtained to assess for cancer in the right lung apex pancreas tumor, thoracic duct in the superior mediastinum. The thoracic duct, which is the major lymphatic vessel in the body, passes through the posterior portion of the superior mediastinum, see Figs 3.87 and 3.92. It enters the superior mediastinum inferiorly, slightly to the left of the midline, having moved to this position just before leaving the posterior mediastinum opposite vertebral level TIV, and continues through the superior mediastinum posterior to the arch of the aorta and the initial portion of the left subclavian artery between the esophagus and the left mediastinal part of the parietal pleura. Posterior mediastinum. The posterior mediastinum is posterior to the pericardial sac and diaphragm and anterior to the bodies of the mid and lower thoracic vertebrae. See figure 3.57. Its superior boundary is a transverse plane passing from the sternal angle to the intervertebral disc between vertebrae TIV and TV. Its inferior boundary is the diaphragm. Laterally, it is bordered by the mediastinal part of parietal pleura on either side. Superiorly, it is continuous with the superior mediastinum. Major structures include in the posterior mediastinum, an esophagus and its associated nerve plexus, and thoracic aorta and its branches, a zygosystem of veins, and a thoracic duct and associated lymph nodes, and sympathetic trunks, and thoracic splanchnic nerves. Esophagus. The esophagus is a muscular tube passing between the pharynx in the neck and the stomach in the abdomen. It begins at the inferior border of the cricoid cartilage, opposite vertebra CVI, and ends at the cardiac opening of the stomach, opposite vertebra TE. The esophagus descends on the anterior aspect of the bodies of the vertebrae, generally in a midline position as it moves through the thorax, figure 3.7. As it approaches the diaphragm, it moves anteriorly and to the left, crossing from the right side of the thoracic aorta to eventually assume a position anterior to it. It then passes through the esophageal hiatus, an opening in the muscular part of the diaphragm at vertebral level TX. The esophagus has a slight anterior to posterior curvature that parallels the thoracic portion of the vertebral column and is secured superiorly by its attachment to the pharynx and inferiorly by its attachment to the diaphragm. Relationships to important structures in the posterior mediastinum. In the posterior mediastinum, the esophagus is related to a number of important structures. The right side is covered by the mediastinal part of the parietal pleura. Posterior to the esophagus, the thoracic duct is on the right side inferiorly, but crosses to the left more superiorly. Also on the left side of the esophagus is the thoracic aorta. Anterior to the esophagus, below the level of the tracheal bifurcation, are the right pulmonary artery and the left main bronchus. The esophagus then passes immediately posteriorly to the left atrium, separated from it only by pericardium. Inferior to the left atrium, the esophagus is related to the diaphragm. Structures other than the thoracic duct posterior to the esophagus include portions of the hemiazygos veins, the right posterior intercostal vessels, and, near the diaphragm, the thoracic aorta. The esophagus is a flexible muscular tube that can be compressed or narrowed by surrounding structures at 4 locations, figure 3.98, the junction of the esophagus with the pharynx and the neck, in the superior mediastinum, where the esophagus is crossed by the arch of the aorta, In the posterior mediastinum, where the esophagus is compressed by the left main bronchus, in the posterior mediastinum, at the esophageal hiatus in the diaphragm. These constrictions have important clinical consequences. For example, a swallowed object is most likely to lodge at a constricted area. An ingested corrosive substance would move more slowly through a narrowed region, causing more damage at this site than elsewhere along the esophagus. Also, constrictions present problems during the passage of medical instruments. Arterial supply and venous and lymphatic drainage. The arterial supply and venous drainage of the esophagus and the posterior mediastinum involve many vessels. Esophageal arteries arise from the thoracic aorta, bronchial arteries, and ascending branches of the left gastric artery in the abdomen. Figure 3.97. Venous drainage involves small vessels returning to the azygos vein, hemiazygos vein, and esophageal branches to the left gastric vein in the abdomen. Lymphatic drainage of the esophagus and the posterior mediastinum returns to posterior mediastinal and left gastric nodes. Innervation. Innervation of the esophagus in general is complex. Esophageal branches arise from the vagus nerves and sympathetic trunks. Striated muscle fibers in the superior portion of the esophagus originate from the branchial arches and are innervated by branchial efferents from the vagus nerves. Smooth muscle fibers are innervated by cranial components of the parasympathetic part of the autonomic division of the peripheral nervous system. Visceral efferents from the vagus nerves. These are preganglionic fibers that synapse in the myenteric and submucosal plexuses of the enteric nervous system in the esophageal wall. Sensory innervation of the esophagus involves visceral afferent fibers originating in the vagus nerves, sympathetic trunks, and splanchnic nerves. The visceral afferents from the vagus nerves are involved in relaying information back to the central nervous system about normal physiological processes and reflex activities. They are not involved in the relay of pain recognition. Figure 3.9. 8 sites of normal esophageal constrictions. The visceral afferents that pass through the sympathetic trunks and the splanchnic nerves are the primary participants in detection of esophageal pain and transmission of this information to various levels of the central nervous system, esophageal plexus. After passing posteriorly to the root of the lungs, the right and left vagus nerves approach the esophagus. As they reach the esophagus, each nerve divides into several branches that spread over this structure, forming the esophageal plexus, figure 3.9. There is some mixing of fibers from the two vagus nerves. As the plexus continues inferiorly on the esophagus toward the diaphragm, just above the diaphragm, fibers of the plexus converge to form two trunks, figure 3.99, esophageal plexus. The anterior vagal trunk on the anterior surface of the esophagus, mainly from fibers originally in the left vagus nerve, turns the posterior vagal trunk on the posterior surface of the esophagus, mainly from fibers originally in the right vagus nerve. The vagal trunks continue on the surface of the esophagus as it passes through the diaphragm into the abdomen. In the clinic, esophageal cancer. When patients present with esophageal cancer, it is important to note which portion of the esophagus contains the tumor, because tumor location determines the sites to which the disease will spread. Figure 3.100. Esophageal cancer spreads quickly to lymphatics, draining to lymph nodes in the neck and around the celiac artery. Endoscopy or barium swallow is used to assess the site. CT and MRI may be necessary to stage the disease. Once the extent of the disease has been assessed, treatment can be planned. In the clinic, esophageal rupture. The first case of esophageal rupture was described by Hermann Boerhaave in 1724. This case was fatal, but early diagnosis has increased the survival rate up to 65%. If the disease is left untreated, mortality is 100%. Treatment is optimal with urgent surgical repair. Typically, the rupture occurs in the lower third of the esophagus, with a sudden rise in intraluminal esophageal pressure produced by vomiting secondary to an uncoordination and failure of the cricopharyngeus muscle to relax. Because the tears typically occur on the left, they are often associated with a large left pleural effusion that contains the gastric contents. In some patients, subcutaneous emphysema may be demonstrated. Thoracic aorta. The thoracic portion of the descending aorta, thoracic aorta, begins at the lower edge of vertebrative, where it is continuous with the arch of the aorta. It ends anterior to the lower edge of vertebratic side, where it passes through the aortic hiatus posterior to the diaphragm. Situated to the left of the vertebral column superiorly, it approaches the midline inferiorly, lying directly anterior to the lower thoracic vertebral body's figure 3.101. Throughout its course, it gives off a number of branches, which are summarized in Table 3.3. Table 3.3 branches of the thoracic aorta: branches, pericardial branches, bronchial branches, esophageal branches, mediastinal branches, posterior intercostal arteries, superior phrenic arteries, subcostal artery, origin and course of few small vessels to the posterior surface of the pericardial sac vary in number, size, and origin. Usually 2 left bronchial arteries from the thoracic aorta and 1 right bronchial artery from the third posterior intercostal artery, or the superior left bronchial artery, 4 or 5 vessels from the anterior aspect of the thoracic aorta, which form a continuous anastomotic chain. Anastomotic connections include esophageal branches of the inferior thyroid artery superiorly and esophageal branches of the left inferior phrenic and the left gastric arteries inferiorly, several small branches supplying lymph nodes, vessels, nerves, and areolar tissue, and the posterior mediastinum, usually 9 pairs of vessels branching from the posterior surface of the thoracic aorta, usually supply lower 9 intercostal spaces. First 2 spaces are supplied by the supreme intercostal artery, a branch of the costocervical trunk, small vessels from the lower part of the thoracic aorta, supplying the posterior part of the superior surface of the diaphragm. They anastomose with the musculophrenic and pericardiophrenic arteries, the lowest pair of branches from the thoracic aorta, located inferior to rib 12. Figure 3.101. A zygos system of veins. The azygos system of veins consists of a series of longitudinal vessels on each side of the body that drain blood from the body wall and move it superiorly to empty into the superior vena cava. Blood from some of the thoracic viscera may also enter the system, and there are anastomotic connections with abdominal veins. The longitudinal vessels may or may not be continuous and are connected to each other from side to side at various points throughout their course. Figure 3.102. The azygos system of veins serves as an important anastomotic pathway capable of returning venous blood from the lower part of the body to the heart if the inferior vena cava is blocked. The major veins in the system are the azygos vein on the right and the hemiazygos vein and the accessory hemiazygos vein on the left. There is significant variation in the origin, course, tributaries, anastomoses, and termination of these vessels. Azygos vein. The azygos vein arises opposite vertebrae or lei at the junction between the right ascending lumbar vein and the right subcostal vein, figure 3.102. It may also arise as a direct branch of the inferior vena cava, which is joined by a common trunk from the junction of the right ascending lumbar vein and the right subcostal vein. The azygos vein enters the thorax through the aortic hiatus of the diaphragm, or it enters through or posterior to the right crus of the diaphragm. It ascends through the posterior mediastinum, usually to the right of the thoracic duct. At approximately vertebral level tiv, it arches anteriorly over the root of the right lung to join the superior vena cava before the superior vena cava enters the pericardial sac. Tributaries of the azygos vein include the right superior intercostal vein, a single vessel formed by the junction of the second, third, and fourth intercostal veins. and 5th to 11th right posterior intercostal veins, the hemiazygos vein, the accessory hemiazygos vein, esophageal veins, and mediastinal veins, pericardial veins, and right bronchial veins, hemiazygos vein. The hemiazygos vein, inferior hemiazygos vein, usually arises at the junction between the left ascending lumbar vein and the left subcostal vein, figure 3.102. It may also arise from either of these veins alone and often has a connection to the left renal vein. The hemiazygos vein usually enters the thorax through the left crus of the diaphragm, but may enter through the aortic hiatus. It ascends through the posterior mediastinum on the left side to approximately vertebral level tics. At this point, it crosses the vertebral column posterior to the thoracic aorta, esophagus, and thoracic duct to enter the azygos vein. Tributaries joining the hemiazygos vein include the lowest 4 or 5 left posterior intercostal veins, esophageal veins, and mediastinal veins. Accessory hemiazygos vein. The accessory hemiazygos vein, superior hemiazygos vein, descends on the left side from the superior portion of the posterior mediastinum to approximately vertebral level TVI, figure 3.102. At this point, it crosses the vertebral column to join the azygos vein, or ends in the hemiazygos vein, or has a connection to both veins. Usually, it also has a connection superiorly to the left superior intercostal vein. Vessels that drain into the accessory hemiazygos vein include 4th to 8th left posterior intercostal veins and sometimes the left bronchial veins, thoracic duct, and the posterior mediastinum. The thoracic duct is the principal channel through which lymph from most of the body is returned to the venous system. It begins as a confluence of lymph trunks in the abdomen, sometimes forming a saccular dilation referred to as the cisterna coeli, child cistern, which drains the abdominal viscera and walls, pelvis, perineum, and lower limbs. The thoracic duct extends from vertebrae to the root of the neck. Entering the thorax posterior to the aorta through the aortic hiatus of the diaphragm, the thoracic duct ascends through the posterior mediastinum to the right of midline between thoracic aorta on the left and the azygos vein on the right, figure 3.103. It lies posterior to the diaphragm and the esophagus and anterior to the bodies of the vertebrae. At vertebral level TV, the thoracic duct moves to the left of midline and enters the superior mediastinum. It continues through the superior mediastinum and into the neck. After being joined, in most cases, by the left jugular trunk, which drains the left side of the head and neck, and the left subclavian trunk, which drains the left upper limb, the thoracic duct empties into the junction of the left subclavian and left internal jugular veins. The thoracic duct usually receives the contents from the confluence of lymph trunks in the abdomen, descending thoracic lymph trunks draining the lower 6 or 7 intercostal spaces on both sides, in upper intercostal lymph trunks draining the upper left 5 or 6 intercostal spaces, in inducts from posterior mediastinal nodes, and in inducts from posterior diaphragmatic nodes. Sympathetic trunks. The sympathetic trunks are an important component of the sympathetic part of the autonomic division of the peripheral nervous system and are usually considered a component of the posterior mediastinum as they pass through the thorax. This portion of the sympathetic trunks consists of 2 parallel cords punctuated by 11 or 12 ganglia, figure 3.104. The ganglia are connected to adjacent thoracic spinal nerves by white and gray rami communicantes and are, figure 3.10, 4 thoracic portion of sympathetic trunks, numbered according to the thoracic spinal nerve with which they are associated. In the superior portion of the posterior mediastinum, the trunks are anterior to the neck of the ribs. Inferiorly, they become more medial in position until they lie on the lateral aspect of the vertebral bodies. The sympathetic trunks leave the thorax by passing posterior to the diaphragm under the medial arcuate ligament, or through the crura of the diaphragm. Throughout their course, the trunks are covered by parietal pleura, branches from the ganglia. Two types of medial branches are given off by the ganglia. The first type includes branches from the upper 5 ganglia. The second type includes branches from the lower 7 ganglia. The first type, which includes branches from the upper 5 ganglia, consists mainly of postganglionic sympathetic fibers which supply the various thoracic viscera. These branches are relatively small and also contain visceral afferent fibers. The second type, which includes branches from the lower 7 ganglia, consists mainly of preganglionic sympathetic fibers, which supply the various abdominal and pelvic viscera. These branches are large, also carry visceral afferent fibers, and form the 3 thoracic splanchnic nerves referred to as the greater, lesser, and least splanchnic nerves, figure 3.104. The greater splanchnic nerve on each side usually arises from the 5th to 9th or 10th thoracic ganglia. It descends across the vertebral bodies, moving in a medial direction, passes into the abdomen through the crus of the diaphragm, and ends in the celiac ganglion. The lesser splanchnic nerve usually arises from the 9th and 10th or 10th and 11th thoracic ganglia. It descends across the vertebral bodies, moving in a medial direction, and passes into the abdomen through the crus of the diaphragm to end in the aortocarinal ganglion. The least splanchnic nerve, lowest splanchnic nerve, usually arises from the 12th thoracic ganglion. It descends and passes into the abdomen through the crus of the diaphragm to end in the renal plexus. Surface anatomy. Thorax surface anatomy. The ability to visualize how anatomical structures in the thorax are related to surface features is fundamental to a physical examination. Landmarks on the body's surface can be used to locate deep structures and to assess function by auscultation and percussion. How to count ribs. Knowing how to count ribs is important because different ribs provide palpable landmarks for the positions of deeper structures. To determine the location of specific ribs, palpate the jugular notch at the superior extent of the manubrium of the sternum. Move down the sternum until a ridge is felt. This ridge is the sternal angle, which identifies the articulation between the manubrium of the sternum and the body of the sternum. The costal cartilage of rib 2 articulates with the sternum at this location. Identify rib second, then continue counting the ribs, moving in a downward and lateral direction, figure 3.105. Figure 3.105, anterior view of chest wall with the locations of skeletal structures shown. A. In women, the location of the nipple relative to a specific intercostal space varies depending on the size of the breasts, which may not be symmetrical. B. In men, note the location of the nipple in the 4th intercostal space. Surface anatomy of the breast in women. Although breasts vary in size, they are normally positioned on the thoracic wall between ribs 2 and bisi and overlie the pectoralis major muscles. Each mammary gland extends superlaterally around the lower margin of the pectoralis major muscle and enters the axilla, figure 3.16. This portion of the gland is the axillary tail or axillary process. The positions of the nipple and areola vary relative to the chest wall depending on breast size. Figure 3.106a. Close-up view of nipple and surrounding areola of the breast. B. Lateral view of the chest wall of a woman showing the axillary process of the breast. Visualizing structures at the TIVV vertebral level. The TV vertebral level is a transverse plane that passes through the sternal angle on the anterior chest wall and the intervertebral disc between TIV and TV vertebrae posteriorly. This plane can easily be located because the joint between the manubrium of the sternum and the body of the sternum forms a distinct bony protuberance that can be palpated. At the TIVV level, figure 3.107, wherein the costal cartilage of rib 2 articulates with the sternum, the superior mediastinum is separated from the inferior mediastinum. The ascending aorta ends, and the arch of the aorta begins. the arch of the aorta ends, and the thoracic aorta begins. The trachea bifurcates. Figure 3.107. Anterior view of the chest wall of a man showing the locations of various structures related to the TIV level, visualizing structures in the superior mediastinum. A number of structures in the superior mediastinum in adults can be visualized based on their positions relative to skeletal landmarks that can be palpated through the skin. Figure 3.18. On each side, the internal jugular and subclavian veins join to form the brachiocephalic veins behind the sternal ends of the clavicles near the sternoclavicular joints. The left brachiocephalic vein crosses from left to right behind the manubrium of the sternum. The brachiocephalic veins unite to form the superior vena cava behind the lower border of the costal cartilage of the right first rib. The arch of the aorta begins and ends at the transverse plane between the sternal angle anteriorly and vertebral level tiv posteriorly. The arch may reach as high as the mid-level of the manubrium of the sternum, the skeleton, visualizing the margins of the heart. Surface landmarks can be palpated to visualize the outline of the heart. Figure 3.109. The upper limit of the heart reaches as high as the third costal cartilage on the right side of the sternum and the second intercostal space on the left side of the sternum. The right margin of the heart extends from the right third costal cartilage to near the right sixth costal cartilage. The left margin of the heart descends laterally from the second intercostal space to the apex, located near the mid-clavicular line in the fifth intercostal space. The lower margin of the heart extends from the sternal end of the right sixth costal cartilage to the apex in the fifth intercostal space near the mid-clavicular line. Where to listen for heart sounds. To listen for valve sounds, position the stethoscope downstream from the flow of blood through the valves. Figure 3.110. The tricuspid valve is heard just to the left of the lower part of the sternum near the fifth intercostal space. The mitral valve is heard over the apex of the heart in the left fifth intercostal space at the mid-clavicular line. And the pulmonary valve is heard over the medial end of the left second intercostal space. And an aortic valve is heard over the medial end of the right second intercostal space. Visualizing the pleural cavities in lungs, pleural recesses, and lung lobes and fissures, palpable surface landmarks can be used to visualize the normal outlines of the pleural cavities and the lungs, and to determine the positions of the pulmonary lobes and fissures. Superiorly, the parietal pleura projects above the first costal cartilage. Anteriorly, the costal pleura approaches the midline posterior to the upper portion of the sternum. Posterior to the lower portion of the sternum, the left parietal pleura does not come as close to the midline as it does on the right side. This is because the heart bulges onto the left side, figure 3.111a. Inferiorly, the pleura reflects onto the diaphragm above the costal margin and courses around the thoracic wall, following in 7XY. Contour, i.e. rib 7th in the mid-clavicular line, rib X in the mid-axillary line, and vertebra TXII posteriorly. The lungs do not completely fill the area surrounded by the pleural cavities, particularly anteriorly and inferiorly. When costomediastinal recesses occur anteriorly, particularly on the left side in relationship to the heart bulge. Costo-diaphragmatic recesses occur inferiorly between the lower lung margin and the lower margin of the pleural cavity. Figure 3.110. Anterior view of the chest wall of a man showing skeletal structures, heart, location of the heart valves, and auscultation points. Figure 3.1. One views of the chest wall showing the surface projections of the lobes and the fissures of the lungs. A. Anterior view in a woman. On the right side, the superior, middle, and inferior lobes are illustrated. On the left side, the superior and inferior lobes are illustrated. B. Posterior view in a woman. On both sides, the superior and inferior lobes are illustrated. The middle lobe on the right side is not visible in this view. In quiet respiration, the inferior margin of the lungs travels around the thoracic wall following a VCC-7 X contour, i.e. rib 6 in the midclavicular line, rib 7 in the midaxillary line, and vertebra TX posteriorly. In the posterior view, the oblique fissure on both sides is located in the midline near the spine of vertebra tiv figs. 3.111 billions and 3.112A. It moves laterally in a downward direction, crossing the 4th and 5th intercostal spaces and reaches rib 6 laterally. In the anterior view, the horizontal fissure on the right side follows the contour of rib 4 and its costal cartilage, and the oblique fissures on both sides follow the contour of rib 6 and its costal cartilage, figure 3.112b. Where to listen for lung sounds. The stethoscope placements for listening for lung sounds are shown in figure 3.113. Figure 3.11, two views of the chest wall. A posterior view in a woman with arms abducted and hands positioned behind her head. On both sides, the superior and inferior lobes of the lungs are illustrated. When the scapula is rotated into this position, the medial border of the scapula parallels the position of the oblique fissure and can be used as a guide for determining the surface projection of the superior and inferior lobes of the lungs. B. Lateral view in a man with his right arm abducted. The superior, middle, and inferior lobes of the right lung are illustrated. The oblique fissure begins posteriorly at the level of the spine of vertebra tiv, passes inferiorly crossing rib 4, the 4th intercostal space, and rib 5th. It crosses the 5th intercostal space at the midaxillary line and continues anteriorly along the contour of rib 6. The horizontal fissure crosses rib V in the midaxillary space and continues anteriorly, crossing the 4th intercostal space and following the contour of rib 4 and its costal cartilage to the sternum, figure 3.1. 1-3 views of the chest wall of a man with stethoscope placements for listening to the lobes of the lungs. A. Anterior views. B. Posterior views. Clinical cases. Case 1. Myocardial infarction. A 65-year-old man was admitted to the emergency room with severe central chest pain that radiated to the neck and predominantly to the left arm. He was overweight and a known heavy smoker. On examination, he appeared gray and sweaty. His blood pressure was 74/40ths, Hg normal range 120/80ths, mmHg. An electrocardiogram ECG was performed and demonstrated anterior myocardial infarction. An urgent echocardiograph demonstrated poor left ventricular function. The cardiac angiogram revealed an occluded vessel, figure 3.114AB. Another approach to evaluating coronary arteries in patients is to perform maximum intensity projection MPCT studies, figure 3.115AB. This patient underwent an emergency coronary artery bypass graft and made an excellent recovery. He has now lost weight, stopped smoking, and exercises regularly. When cardiac cells die during a myocardial infarction, pain fibers, visceral afferents, are stimulated. These visceral sensory fibers follow the course of sympathetic fibers that innervate the heart and enter the spinal cord between the TI and TIV levels. At this level, somatic afferent nerves from spinal nerves T1 to T4 also enter the spinal cord via the posterior roots. Both types of afferents, visceral and somatic, synapse with inner neurons, which then synapse with second neurons whose fibers pass across the cord and then ascend to the somatosensory areas of the brain that represent the T1 to T4 levels. The brain is unable to distinguish clearly between the visceral sensory distribution and the somatic sensory distribution, and therefore the pain is interpreted as arising from the somatic regions rather than the visceral organ, i.e. the heart, figure 3.114C. The patient was breathless because his left ventricular function was poor. When the left ventricle fails, it produces two effects. First, the contractile force is reduced. This reduces the pressure of the ejected blood and lowers the blood pressure. The left atrium has to work harder to fill the failing left ventricle. This extra work increases left atrial pressure, which is reflected in increased pressure in the pulmonary veins, and this subsequently creates a higher, figure 3.114, A. Normal left coronary artery angiogram, B. Left coronary artery angiogram showing decreased flow due to blockages. Case 1 conted, figure 3.114, Conce mechanism for perceiving heart pain in tone to 4 dermatones, pulmonary venular pressure. This rising pressure will cause fluid to leak from the capillaries into the pulmonary interstitium and then into the alveoli. Such fluid is called pulmonary edema, and it markedly restricts gas exchange. This results in shortness of breath. This man had a blocked left coronary artery, as shown in Fig. 3.114 billions. It is important to know which coronary artery is blocked. The left coronary artery supplies the majority of the left side of the heart. The left main stem vessel is approximately 2 centimeters long and divides into the circumflex artery, which lies between the atrium and the ventricle, in the coronary sulcus, and the anterior interventricular artery, which is often referred to as the left anterior descending artery LAD. When the right coronary artery is involved with arterial disease and occludes, associated disorders of cardiac rhythm often result because the sinuatrial and the atrioventricular nodes derive their blood supplies predominantly from the right coronary artery. When this patient sought medical care, his myocardial function was assessed using ECG, echocardiography, and angiography. During a patient's initial examination, the physician will usually assess myocardial function. After obtaining a clinical history and carrying out a physical examination, a differential diagnosis for the cause of the malfunctioning heart is made. Objective assessment of myocardial and valve function is obtained in the following ways. ECG electrocardiography, a series of electrical traces taken around the long and short axes of the heart that reveal heart rate and rhythm and conduction defects. In addition, it demonstrates the overall function of the right and left sides of the heart and points of dysfunction. Specific changes in the ECG relate to the areas of the heart that have been involved in a myocardial infarction. For example, a right coronary artery occlusion produces infarction in the area of myocardium it supplies, which continues. Case 1 Kant is predominantly the inferior aspect. The infarct is therefore called an inferior myocardial infarction. The ECG changes are demonstrated in the leads that visualize the inferior aspect of the myocardium, namely leads 2, and AVF. Chest radiography reveals the size of the heart and chamber enlargement. Careful observation of the lungs will demonstrate excess fluid pulmonary edema, which builds up when the left ventricle fails and can produce marked respiratory compromise and death unless promptly treated. In blood tests, the heart releases enzymes during myocardial infarction, namely lactate dehydrogenase LDH, creatine kinase CK, and aspartate transaminase OSTAT. These plasma enzymes are easily measured in the hospital laboratory and used to determine the diagnosis at an early stage. Further specific enzymes termed isoenzymes can also be determined. Creatine kinase MB, isoenzyme CKMB. Radiography reveals the size of the heart. The ECG changes are demonstrated in the leads that visualize the inferior aspect of the myocardium, namely leads 2, and AVF. Chest radiography reveals the size of the heart and chamber enlargement. Careful observation of the lungs will demonstrate excess fluid pulmonary edema, which builds up when the left ventricle fails and can produce marked respiratory compromise and death unless promptly treated. When blood tests, the heart releases enzymes during myocardial infarction, namely lactate dehydrogenase LDH, creatine kinase CK, and aspartate transaminase AST. These plasma enzymes are easily measured in the hospital laboratory and used to determine the diagnosis at an early stage. Further specific enzymes, termed isoenzymes, can also be determined. Creatine kinase MB isoenzyme, CKMB. Newer tests include an assessment for troponin, a specific component of the myocardium which is released when cardiac cells die during myocardial infarction. Exercise testing. Patients are connected to an ECG monitor and exercised on a treadmill. Areas of ischemia or poor blood flow can be demonstrated, so localizing the vascular abnormality. Nuclear medicine. Thallium, a radioactive X-ray emitter, and its derivatives are potassium analogs. They are used to determine areas of coronary ischemia. If no areas of myocardial uptake are demonstrated when these substances are administered to a patient, the myocardium is dead. Coronary angiography. Small arterial catheters are maneuvered from a femoral artery puncture site through the femoral artery and aorta and up to the origins of the coronary vessels. X-ray contrast medium is then injected to demonstrate the coronary vessels and their important branches. If there is any narrowing stenosis, angioplasty may be carried out. In angioplasty, tiny balloons are passed across the narrowed areas and inflated to refashion the vessel and so prevent further coronary ischemia and myocardial infarction. Figure 3.115. Axial maximum intensity projection MBT image through the heart. A. Normal anterior interventricular left anterior descending artery. B. Stenotic calcified anterior interventricular left anterior descending artery. Case 2. Pulmonary embolism. A 53-year-old man presented to the emergency department with a 5-hour history of sharp pleuritic chest pain and shortness of breath. The day before, he was on a long-haul flight, returning from his holidays. He was usually fit and well and was a keen mountain climber. He had no previous significant medical history. On physical examination, his lungs were clear. He was tachypneic at 24 min, and his saturation was reduced to 92% on room air. Pulmonary embolism was suspected, and the patient was referred for a CT pulmonary angiogram. The study demonstrated clots within the right and left main pulmonary arteries. There was no pleural effusion, lung collapse, or consolidation. He was immediately started on subcutaneous enoxaparin and converted to oral anticoagulation over the course of a couple of days. The whole treatment lasted 6 months as no other risk factors except immobilization during a long-haul flight were identified. There were no permanent sequelae. The embolic material usually originates in the peripheral deep veins of the lower limbs and less commonly in the pelvic, renal, or upper limb deep veins. The material gets detached from the main thrombus in the deep veins and travels into the pulmonary circulation, where it can lodge either in the pulmonary trunk and main pulmonary arteries, giving rise to central pulmonary embolism, or in the lobar, segmental, or subsegmental branches, giving rise to peripheral embolism. The gravity of symptoms is partly dependent on the thrombus load and on which part of the pulmonary arterial tree is affected. Large pulmonary embolisms can lead to severe hemodynamic and respiratory compromise and death, e.g., a saddle thrombus lodged in the pulmonary trunk and in both main pulmonary arteries. Common risk factors include immobilization, surgery, trauma, malignancy, pregnancy, oral contraceptives, and hereditary factors. Case 3. Cervical rib. A young man has black areas of skin on the tips of his fingers of his left hand. A clinical diagnosis of platelet emboli was made and a source of the emboli sought. Emboli can arise from many sources. There are clots and plugs of tissue, usually platelets, that are carried from a source to eventually reside in small vessels which they may occlude. Arterial emboli may arise in the heart or in the arteries that supply the region affected. In cases of infected emboli, bacteria grow on the valve and are showered off into the peripheral circulation. A neck radiograph and coronal CT image of the neck demonstrates a cervical rib. Figure 3 may produce 3 distinct disease entities. In arterial compression and embolization, the cervical rib or band on the undersurface of the distal portion of the subclavian artery reduces the diameter of the vessel and allows eddy currents to form. Platelets aggregate and atheroma may develop in this region. This debris can be dislodged and flow distally within the upper limb vessels to block off blood flow to the fingers and the hand, a condition called distal embolization, tension on the T1 nerve. The T1 nerve, which normally passes over rib Y, is also elevated by the presence of a cervical rib. Thus, the patient may experience a sensory disturbance over the medial aspect of the forearm and develop wasting of the intrinsic muscles of the hand. Compression of the subclavian vein. This may induce axillary vein thrombosis. A Doppler ultrasound scan revealed marked stenosis of the subclavian artery at the outer border of the rib with abnormal flow distal to the narrowing. Within this region of abnormal flow, there was evidence of thrombus adherent to the vessel wall. This patient underwent surgical excision of the cervical rib and had no further symptoms. A figure 3.116 cervical ribs. A neck radiograph demonstrating bilateral cervical ribs. B coronal computed tomography image showing cervical ribs. Case 4. Lung cancer. A 52-year-old man presented with headaches and shortness of breath. He also complained of coughing up small volumes of blood. Clinical examination revealed multiple dilated veins around the neck. A chest radiograph demonstrated an elevated diaphragm on the right and a tumor mass, which was believed to be a primary bronchogenic carcinoma. By observing the clinical findings and applying anatomical knowledge, the site of the tumor can be inferred. Case 5. Chest wound. A 35-year-old man was shot during an armed robbery. The bullet entry wound was in the right fourth intercostal space above the nipple. A chest radiograph obtained on admission to the emergency room demonstrated complete collapse of the lung. A further chest radiograph performed 20 minutes later demonstrated an air fluid level in the pleural cavity, a figure 3.117, EFIG. 3.117 chest radiograph demonstrating an air fluid level in the pleural cavity. The multiple dilated veins around the neck are indicative of venous obstruction. The veins are dilated on both sides of the neck, implying that the obstruction must be within a common vessel, the superior vena cava. Anterior to the superior vena cava in the right side of the chest is the phrenic nerve, which supplies the diaphragm. Because the diaphragm is elevated, suggesting paralysis, it is clear that the phrenic nerve has been involved with the tumor. 3 common pathological processes may occur in the pleural cavity if air is introduced into the pleural cavity. A pneumothorax develops and the lung collapses because of its own elastic recoil. The pleural space fills with air, which may further compress the lung. Most patients with a collapsed lung are unlikely to have respiratory impairment. Under certain conditions, air may enter the pleural cavity at such a rate that it shifts and pushes the mediastinum to the opposite side of the chest. This is called tension pneumothorax and is potentially lethal, requiring urgent treatment by insertion of an intercostal tube to remove the air. The commonest causes of pneumothorax are rib fractures and positive pressure ventilation lung damage. The pleural cavity may fill with fluid of pleural effusion, and this can be associated with many diseases, e.g. lung infection, cancer, abdominal sepsis. It is important to aspirate fluid from these patients to relieve any respiratory impairment and to carry out laboratory tests on the fluid to determine its nature. Severe chest trauma can lead to development of hemopneumothorax. A tube must be inserted to remove the blood and air that has entered the pleural space and prevent respiratory impairment. This man needs treatment to drain either the air or fluid or both. The pleural space can be accessed by passing a needle between the ribs into the pleural cavity. In a normal, healthy adult, the pleural space is virtually non-existent. Therefore, any attempt to introduce a needle into this space is unlikely. Case 5, Kant. To succeed in the procedure may damage the underlying lung. Before any form of chest tube is inserted, the rib must be well anesthetized by infiltration because its periosteum is extremely sensitive. The intercostal drain should pass directly on top of the rib. Insertion adjacent to the lower part of the rib may damage the artery, vein, and nerve, which lie within the neurovascular bundle. Appropriate sites for insertion of a chest drain are either in the fourth or fifth intercostal space between the anterior axillary and mid-axillary anatomical lines. This position is determined by palpating the sternal angle, which is the point of articulation of rib second counting. Inferiorly will determine the rib number, and simple observation will determine the positions of the anterior axillary and mid-axillary lines. Insertion of any tube or needle below the fifth interspace runs an appreciable risk of crossing the pleural recesses and placing the needle or the drain into either the liver or the spleen, depending upon which side the needle is inserted. Case 6. Broken pacemaker. An elderly woman was admitted to the emergency room with severe cardiac failure. She had a left-sided pacemaker box, which had been inserted for a cardiac rhythm disorder, fast atrial fibrillation, many years previously. An ECG demonstrated fast atrial fibrillation. A chest radiograph showed that the wire from the pacemaker had broken under the clavicle. Anatomical knowledge of this region of the chest explains why the wire broke. Many patients have cardiac pacemakers. A wire rises from the pacemaker, which lies within the subcutaneous tissue over the pectoralis major muscle, and travels from the pacemaker under the skin to pierce the axillary vein, just beneath the clavicle, lateral to the subclavius muscle. The wire then passes through the subclavian vein, the brachiocephalic vein, the superior vena cava, and the right atrium, and lies on the wall of the right ventricle, where it can stimulate the heart to contract, a figure 3.18. If the wire pierces the axillary vein directly adjacent to the subclavius muscle, it is possible that after many years of shoulder movement, the subclavius muscle stresses and breaks the wire, causing the pacemaker to fail. Every effort is made to place the insertion point of the wire as far laterally as feasible within the first part of the axillary vein. A figure 3.118 chest radiograph of an individual with a pacemaker. The pacemaker wires, too, can be seen traveling through the venous system to the heart, where one ends in the right atrium and the other ends in the right ventricle. Case 7. Coarctation of the aorta. A 20-year-old man visited his family doctor because he had a cough. A chest radiograph demonstrated translucent notches along the inferior border of ribs 2 to vice, a figure 3.119. He was referred to a cardiologist, and a diagnosis of coarctation of the aorta was made. The rib notching was caused by dilated collateral intercostal arteries. Coarctation of the aorta is a narrowing of the aorta distal to the left subclavian artery. This narrowing can markedly reduce blood flow to the lower body. Many of the vessels above the narrowing therefore enlarge due to the increased pressure so that blood can reach the aorta below the level of the narrowing. Commonly, the internal thoracic, superior, epigastric, and musculophrenic arteries enlarge anteriorly. These arteries supply the anterior intercostal arteries, which anastomose with the posterior intercostal arteries that allow blood to flow retrogradely into the aorta. Enlargement of the intercostal vessels results in notching of the ribs. The first and second posterior intercostal vessels are supplied from the costocervical trunk, which arises from the subclavian artery proximal to the coarctation, so do not enlarge and do not induce rib notching. EFIG 3.19. Chest radiograph demonstrating translucent notches along the inferior border of ribs 2 to 6, case 8. Aortic dissection. A 62-year-old man was admitted to the emergency room with severe interscapular pain. His past medical history indicated that he was otherwise fit and well. However, it was noted he was 6 feet 9 inches and had undergone previous eye surgery for dislocating lenses. On examination, the man was pale, clammy, and hypotensive. The pulse in his right groin was weak. An ECG demonstrated an inferior myocardial infarction. Serum blood tests revealed poor kidney function and marked acidosis. The patient was transferred to the CT scanner, and a diagnosis of aortic dissection was made. Aortic dissection is an uncommon disorder in which a small tear occurs within the aortic wall, a figure 3.120. The aortic wall contains 3 layers: an intima, a media, and an adventitia. A tear in the intima extends into the media and peels it away, forming a channel within the wall of the vessel. Usually the blood re-enters the main vessel wall distal to its point of entry. The myocardial infarction. Aortic dissection may extend retrogradely to involve the coronary sinus of the right coronary artery. Unfortunately, in this patient's case, the right coronary artery became occluded as the dissection passed into the origin. In normal individuals, the right coronary artery supplies the anterior-inferior aspect of the myocardium, and this is evident as an anterior myocardial infarct on an ECG. The ischemic left leg. The 2 channels within the aorta have extended throughout the length of the aorta into the right iliac system and to the level of the right femoral artery. Although blood flows through these structures, it often causes reduced blood. Case 8. Cont. Flow. Hence, the reduced blood flow into the left lower limb renders it ischemic. The patient became acidotic. All cells in the body produce acid, which is excreted in the urine or converted into water with the production of carbon dioxide, which is removed with ventilation. Unfortunately, when organs become extremely ischemic, they release significant amounts of hydrogen ions. Typically, this occurs when the gut becomes ischemic. With the pattern of dissection, 1. The celiac trunk, superior mesenteric artery, and inferior mesenteric artery can be effectively removed from the circulation, or 2. The blood flow within these vessels can be significantly impeded, rendering the gut ischemic and hence accounting for the relatively high hydrogen ion levels. Kidney ischemia. Similarly, the dissection can impair blood flow to the kidneys, which decreases their ability to function. Treatment. The patient underwent emergency surgery and survived. Interestingly, the height of the patient and the previous lens surgery would suggest a diagnosis of Marfan syndrome, and a series of blood tests and review of the family history revealed this was so. EFIG 3.120. A. CT image of aortic dissection. B. Normal aorta left and an aortic dissection right. The line in the right figure indicates the plane of the CT scan shown in A. Case 9. Pneumonia. A 35-year-old male patient presented to his family practitioner because of recent weight loss, 14 lb, over the previous 2 months. He also complained of a cough with streaks of blood in the sputum hemoptysis and left-sided chest pain. Recently, he noticed significant sweating, especially at night, which necessitated changing his sheets. On examination, the patient had a low-grade temperature and was tachypnic, breathing fast. There was reduced expansion of the left side of the chest. When the chest was percussed, it was noted that the anterior aspect of the left chest was dull compared to the resonant percussion note of the remainder of the chest. Auscultation listening with a stethoscope revealed decreased breath sounds, which were hoarse in nature, bronchial breathing. A diagnosis of chest infection was made. Chest infection is a common disease. In most patients, the infection affects the large airways and bronchi. If the infection continues, exudates and transudates are produced, filling the alveoli and the secondary pulmonary lobules. The diffuse patchy nature of this type of infection is termed bronchial pneumonia. Given the patient's specific clinical findings, bronchial pneumonia was unlikely. From the clinical findings, it was clear that the patient was likely to have a pneumonia confined to a lobe. Because there are only 2 lobes in the left lung, the likely diagnosis was a left upper lobe pneumonia. A chest radiograph was obtained, a figure 3.121. The posterior-anterior view of the chest demonstrated an area of veil-like opacification throughout the whole of the left lung. Knowing the position of the oblique fissure, any consolidation within the left upper lobe will produce this. Veil-like shadowing, lateral radiographs are usually not necessary, but would demonstrate opacification anteriorly and superiorly that ends abruptly at the oblique fissure. Upper lobe pneumonias are unusual because most patients develop gravity-dependent infection. Certain infections, however, are typical within the middle and upper lobes, commonly tuberculosis, TB, and histoplasmosis. A review of the patient's history suggested a serious and chronic illness, and the patient was admitted to hospital. After admission, a bronchoscopy was carried out, and sputum was aspirated from the left upper lobe bronchus. This was cultured in the laboratory and also viewed under the microscope, and tuberculous bacilli TB were identified. A figure 3.12 one-chest radiograph showing left upper lobe infection. Case 10, esophageal cancer. A 68-year-old man came to his family physician complaining of discomfort when swallowing, dysphagia. The physician examined the patient and noted since his last visit, he had lost approximately 18 lb over 6 months. Routine blood tests revealed the patient was anemic, and he was referred to the gastroenterology unit. A diagnosis of esophageal cancer was made, and the patient underwent a resection, which involved a chest and abdominal incision. After 4 years, the patient remains well, though still subject to follow-up. The patient underwent a flexible endoscopic examination of the esophagus, in which a tube is placed through the mouth and into the esophagus, and a camera is placed on the end of the tube. It is also possible to use biopsy forceps to obtain small portions of tissue for adequate diagnosis. Diagnosis of esophageal carcinoma was made squamous cell type, and the patient underwent a staging procedure. Staging of any malignancy is important because it determines the extent of treatment and allows the physician to determine the patient's prognosis. In this case, our patient underwent a CT scan of the chest and abdomen, which revealed no significant lymph nodes around the lower third esophageal tumor. The abdominal scan revealed no evidence of spread to the nodes around the celiac trunk and no evidence of spread to the liver. Bleeding was the cause of the anemia. Many tumors of the gastrointestinal system are remarkably friable, and with the passage of digested material across the tumor, low-grade chronic bleeding occurs. Over a period of time, the patient is rendered anemic, which in the first instance is asymptomatic. However, it can be diagnosed on routine blood tests. Complex surgery is planned. The length of the esophagus is approximately 22 centimeters. Tumor spread can occur through the submucosal route and also through locoregional lymph nodes. The lymph nodes drain along the arterial supply to the esophagus, which is predominantly supplied by the inferior thyroid artery. Esophageal branches from the thoracic aorta and branches from the left gastric artery. The transthoracic esophagectomy procedure involves placing the patient supine. A laparotomy is performed to assess for any evidence of disease in the abdominal cavity. The stomach is mobilized. With preservation of the right gastric and right gastromental arteries, the short gastric vessels and left gastric vessels are divided, and a pyloromyotomy is also performed. The abdominal wound is then closed, and the patient is placed in the left lateral position. A right posterolateral thoracotomy is performed through the fifth intercostal space, and the azygos vein is divided to provide full access to the whole length of the esophagus. The stomach is delivered through the diaphragmatic hiatus. The esophagus is resected, and the stomach is anastomosed to the cervical esophagus. The patient made an uneventful recovery. Most esophageal cancers are diagnosed relatively late and often have lymph node metastatic spread. A number of patients will also have a spread of tumor to the liver. The overall prognosis for esophageal cancer is poor, with approximately a 25% 5-year survival rate. Diagnosing esophageal cancer in its early stages before lymph node spread is ideal and can produce a curative procedure. Our patient went on to have chemotherapy and enjoys a good quality of life 4 years after his operation. Case 11, venous access. A 45-year-old woman with a history of breast cancer in the left breast returned to her physician. Unfortunately, the disease had spread to the axillary lymph nodes and bones, bony metastatic disease. A surgeon duly resected the primary breast tumor with a wide local excision and then performed an axillary nodal clearance. The patient was then referred to an oncologist for chemotherapy. Chemotherapy was delivered through a portacath, which is a subcutaneous reservoir from which a small catheter passes under the skin into the internal jugular vein. The patient duly underwent a portacath insertion without complication, completed her course of chemotherapy, and is currently doing well 5 years later. The portacath was placed on the patient's right anterior chest wall, and the line was placed into the right internal jugular vein. The left internal jugular vein and subcutaneous tissues were not used. The reason for not using this site was that the patient had previously undergone an axillary dissection on the left, and the lymph nodes and lymphatics were removed. Placement of a portacath in this region may produce an inflammatory response and may even get infected. Unfortunately, because there are no lymphatics to drain away infected material and to remove bacteria, severe sepsis and life-threatening infection may ensue. How was it placed? The ultrasound shows an axial image across the root of the neck on the right, demonstrating the right common carotid. Case 12, cystic fibrosis with bronchiectasis. A 15-year-old girl presented to the emergency department with a 1-week history of productive cough with copious purulent sputum, increasing shortness of breath, fatigue, fever around 38.5 degrees Celsius, and no response to oral amoxicillin prescribed to her by a family physician. The patient was diagnosed with cystic fibrosis shortly after birth and had multiple admissions to the hospital for pulmonary and gastrointestinal manifestations of the disease. Physical examination on the current admission to the ER revealed widespread inspiratory crackles, mild tachycardia of 105 min, and fever of 38.2 degrees Celsius. Diagnosis of infective exacerbation of bronchiectasis was made. Sputum was sent for microbiology, which later came back positive for Pseudomonas aeruginosa, a common pathogen isolated in such patients. Cystic fibrosis is an autosomal recessive disorder affecting the function of exocrine glands due to a gene mutation, leading to an abnormally low concentration of chloride in artery in the right internal jugular vein. The internal jugular vein is the larger of the two structures and generally demonstrates normal respiratory variation, compressibility, and a size dependence upon the patient's position. When the patient is placed in the head-down position, the vein fills and makes puncture easy. The risks of the procedure. As with all procedures and operations, there is always a small risk of complication. These risks are always balanced against the potential benefits of the procedure. Placing the needle into the internal jugular vein can be performed under ultrasound guidance, which reduces the risk of puncturing the common carotid artery. Furthermore, by puncturing under direct vision, it is less likely that the operator will hit the lung apex and pierce the superior pleural fascia, which may produce a pneumothorax. The position of the indwelling catheter. The catheter is placed through the right internal jugular vein and into the right brachiocephalic vein. The tip of the catheter is then placed more inferiorly at the junction of the right atrium and the superior vena cava. The reason for placing the catheter in such a position relates to the agents that are infused. Most chemotherapeutic agents are severely cytotoxic kill cells, and enabling good mixing with the blood prevents thrombosis and vein wall irritation. Exocrine secretions, rendering them thick and sticky. Thick secretions cause blockage and subsequent damage to the airways, bowel, pancreas, liver, and reproductive tract. In the lungs, thick non-clearing secretions lead to recurrent infections and persistent inflammation, resulting in permanent distortion and dilation of the distal bronchi, a condition known as bronchiectasis. Bronchiectasis can be seen on plain chest radiographs as tubular tram track-like structures, particularly affecting the upper lobes. Computed tomography can easily demonstrate the extent of airway damage and identify potential pulmonary complications of cystic fibrosis, such as lobar collapse, pneumothorax, or enlargement of the pulmonary trunk due to pulmonary hypertension. The patient was admitted for a course of broad-spectrum intravenous antibiotics and intensive chest physiotherapy, and made satisfactory recovery from the acute episode. She was discharged home on oral prophylactic antibiotics with an ongoing physiotherapy program. Conceptual overview. General description. The abdomen is a roughly cylindrical chamber extending from the inferior margin of the thorax to the superior margin of the pelvis and the lower limb. Figure 4.1a. The inferior thoracic aperture forms a superior opening to the abdomen and is closed by the diaphragm. Inferiorly, the deep abdominal wall is continuous with the pelvic wall at the pelvic inlet. Superficially, the inferior limit of the abdominal wall is the superior margin of the lower limb. The chamber enclosed by the abdominal wall contains a single large peritoneal cavity, which freely communicates with the pelvic cavity. Figure 4.1 Abdomen. A. Boundaries. Abdominal viscera are either suspended in the peritoneal cavity by mesenteries or positioned between the cavity and the musculoskeletal wall. Figure 4.1b. Abdominal viscera include on major elements of the gastrointestinal system, the caudal end of the esophagus, stomach, small and large intestines, liver, pancreas, and gallbladder, and the spleen, components of the urinary system, kidneys and ureters, and the suprarenal glands, and major neurovascular structures, functions, houses, and protects major viscera. The abdomen houses major elements of the gastrointestinal system. Figure 4.2, the spleen, and parts of the urinary system. Much of the liver, gallbladder, stomach, and spleen, and parts of the colon are under the domes of the diaphragm, which project superiorly above the costal margin of the thoracic wall, and as a result, these abdominal viscera are protected by the thoracic wall. The superior poles of the kidneys are deep to the lower ribs. Viscera not under the domes of the diaphragm are supported and protected predominantly by the muscular walls of the abdomen. Breathing. One of the most important roles of the abdominal wall is to assist in breathing. It relaxes during inspiration to accommodate expansion of the thoracic cavity and the inferior displacement of abdominal viscera during contraction of the diaphragm, figure 4.3. During expiration, it contracts to assist in elevating the domes of the diaphragm, thus reducing thoracic volume. Material can be expelled from the airway by forced expiration using the abdominal muscles, as in coughing or sneezing. Changes in intra-abdominal pressure. Contraction of abdominal wall muscles can dramatically increase intra-abdominal pressure when the diaphragm is. Figure 4.4. Increasing intra-abdominal pressure to assist in micturition, defecation, and childbirth. In a fixed position, figure 4.4. Air is retained in the lungs by closing valves in the larynx and the neck. Increased intra-abdominal pressure assists in voiding the contents of the bladder and rectum and in giving birth. Component parts. Wall. The abdominal wall consists partly of bone, but mainly of muscle, figure 4.5. The skeletal elements of the wall, figure 4.5a, are the 5 lumbar vertebrae and their intervening intervertebral discs, the superior expanded parts of the pelvic bones, and in bony components of the inferior thoracic wall, including the costal margin, rib swells, the end of rib sheet, and the xiphoid process. Muscles make up the rest of the abdominal wall, figure 4.5b, lateral to the vertebral column. The quadratus lumborum, psoas major, and iliacus muscles reinforce the posterior aspect of the wall. The distal ends of the psoas major and iliacus muscles pass into the thigh and are major flexors of the hip joint. Lateral parts of the abdominal wall are predominantly formed by 3 layers of muscles, which are similar in orientation to the intercostal muscles of the thorax: transversus abdominis, internal oblique, and external oblique. Figure 4.5 Abdominal wall. A. Skeletal elements. B. Muscles. Abdomen. Anteriorly, a segmented muscle, the rectus abdominis, on each side, spans the distance between the inferior thoracic wall and the pelvis. Structural continuity between posterior, lateral, and anterior parts of the abdominal wall is provided by thick fascia posteriorly and by flat tendinous sheets, aponeuroses, derived from muscles of the lateral wall. A fascial layer of varying thickness separates the abdominal wall from the peritoneum, which lines the abdominal cavity. Abdominal cavity. The general organization of the abdominal cavity is one in which a central gut tube gastrointestinal system is suspended from the posterior abdominal wall and partly from the anterior abdominal wall by thin sheets of tissue, mesenteries, figure 4.6, a ventral anterior mesentery for proximal regions of the gut tube, a dorsal posterior mesentery along the entire length of the system. Different parts of these two mesenteries are named according to the organs they suspend or with which they are associated. Major viscera, such as the kidneys, that are not suspended in the abdominal cavity by mesenteries are associated with the abdominal wall. The abdominal cavity is lined by peritoneum, which consists of an epithelial-like single layer of cells, the mesothelium, together with a supportive layer of connective tissue. Peritoneum is similar to the pleura and serous pericardium in the thorax. The peritoneum reflects off the abdominal wall to become a component of the mesenteries that suspend the viscera. And parietal peritoneum lines the abdominal wall. And visceral peritoneum covers suspended organs. Normally, elements of the gastrointestinal tract and its derivatives completely fill the abdominal cavity, making the peritoneal cavity a potential space, and visceral peritoneum on organs and parietal peritoneum on the adjacent abdominal walls slide freely against one another. Abdominal viscera are either intraperitoneal or retroperitoneal. Figure 4.6. The gut tube is suspended by mesenteries, intraperitoneal structures, such as elements of the gastrointestinal system, are suspended from the abdominal wall by mesenteries, and structures that are not suspended in the abdominal cavity by a mesentery and that lie between the parietal peritoneum and abdominal wall are retroperitoneal in position. Retroperitoneal structures include the kidneys and ureters, which develop in the region between the peritoneum and the abdominal wall and remain in this position in the adult. During development, some organs, such as parts of the small and large intestines, are suspended initially in the abdominal cavity by a mesentery and later become retroperitoneal secondarily by fusing with the abdominal wall, figure 4.7, showing the progression A to C from an intraperitoneal organ to A. Large vessels, nerves, and lymphatics are associated with the posterior abdominal wall along the median axis of the body in the region where, during development, the peritoneum reflects off the wall as the dorsal mesentery, which supports the developing gut tube. As a consequence, branches of the neurovascular structures that pass to parts of the gastrointestinal system are unpaired, originate from the interior aspects of their parent structures, and travel in mesenteries or pass retroperitoneally in areas where the mesenteries secondarily fuse to the wall. Generally, vessels, nerves, and lymphatics to the abdominal wall into organs that originate as retroperitoneal structures branch laterally from the central neurovascular structures and are usually paired, one on each side. Inferior thoracic aperture. The superior aperture of the abdomen is the inferior thoracic aperture, which is closed by the diaphragm CPP 126 to 127. The margin of the inferior thoracic aperture consists of vertebra texiad, ribs poive, the distal end of rib sheath, the costal margin, and the xiphoid process of the sternum. Diaphragm. The musculotendinous diaphragm separates the abdomen from the thorax. The diaphragm attaches to the margin of the inferior thoracic aperture, but the attachment is complex posteriorly and extends into the lumbar area of the vertebral column, figure 4.8. On each side, a muscular extension cruce firmly anchors the diaphragm to the anterolateral surface of the vertebral column as far down as vertebra Lee on the right and vertebra Lee on the left. Because the costal margin is not complete posteriorly, the diaphragm is anchored to arch-shaped arcuate ligaments, which span the distance between available bony points and the intervening soft tissues. And medial and lateral arcuate ligaments cross muscles of the posterior abdominal wall and attach to vertebrae, the transverse processes of vertebrae and ribs sold, respectively. A median arcuate ligament crosses the aorta and is continuous with the crus on each side. The posterior attachment of the diaphragm extends much farther inferiorly than the anterior attachment. Consequently, the diaphragm is an important component of the posterior abdominal wall, to which a number of viscera are related. Pelvic inlet. The abdominal wall is continuous with the pelvic wall at the pelvic inlet, and the abdominal cavity is continuous with the pelvic cavity. The circular margin of the pelvic inlet is formed entirely by bone, and posteriorly by the sacrum, unanteriorly by the pubic symphysis, and laterally on each side by a distinct bony rim on the pelvic bone, figure 4.9. Because of the way in which the sacrum and attached pelvic bones are angled posteriorly on the vertebral column, the pelvic cavity is not oriented in the same vertical plane as the abdominal cavity. Instead, the pelvic cavity projects posteriorly, and the inlet opens anteriorly and somewhat superiorly, figure 4.10. Relationship to other regions. Thorax. The abdomen is separated from the thorax by the diaphragm. Structures pass between the two regions through or posterior to the diaphragm. See figure 4.8. Pelvis. The pelvic inlet opens directly into the abdomen, and structures pass between the abdomen and pelvis through it. The peritoneum lining the abdominal cavity is continuous with the peritoneum in the pelvis. Consequently, the abdominal cavity is entirely continuous with the pelvic cavity, figure 4.11. Infections in one region can therefore freely spread into the other. The bladder expands superiorly from the pelvic cavity into the abdominal cavity, and during pregnancy, the uterus expands freely superiorly out of the pelvic cavity into the abdominal cavity. Lower limb. The abdomen communicates directly with the thigh through an aperture formed anteriorly between the inferior margin of the abdominal wall, marked by the inguinal ligament, and the pelvic bone, figure 4.12. Structures that pass through this aperture are a major artery and vein of the lower limb, the femoral nerve, which innervates the quadriceps femoris muscle, which extends the knee, lymphatics, and a distal lens of psoas major and iliacus muscles, which flex the thigh at the hip joint. As vessels pass inferior to the inguinal ligament, their names change. The external iliac artery and vein of the abdomen become the femoral artery and vein of the thigh. Figure 4.1. Two structures passing between the abdomen and thigh. Key features: arrangement of abdominal viscera in the adult. A basic knowledge of the development of the gastrointestinal tract is needed to understand the arrangement of viscera and mesenteries in the abdomen, figure 4.13. The early gastrointestinal tract is oriented longitudinally in the body cavity and is suspended from surrounding walls by a large dorsal mesentery and a much smaller ventral mesentery. Superiorly, the dorsal and ventral mesenteries are anchored to the diaphragm. The primitive gut tube consists of the foregut, the midgut, and the hindgut. Massive longitudinal growth of the gut tube, rotation of selected parts of the tube, and secondary fusion of some viscera and their associated mesenteries to the body wall participate in generating the adult arrangement of abdominal organs. Development of the foregut. In abdominal regions, the foregut gives rise to the distal end of the esophagus, the stomach, and the proximal part of the duodenum. The foregut is the only part of the gut tube suspended from the wall by both the ventral and dorsal mesenteries. A diverticulum from the anterior aspect of the foregut grows into the ventral mesentery, giving rise to the liver and gallbladder, and ultimately to the ventral part of the pancreas. The dorsal part of the pancreas develops from an outgrowth of the foregut into the dorsal mesentery. The spleen develops in the dorsal mesentery in the region between the body wall and presumptive stomach. In the foregut, the developing stomach rotates clockwise and the associated dorsal mesentery containing the spleen moves to the left and greatly expands. During this process, part of the mesentery becomes associated with and secondarily fuses with the left side of the body wall. At the same time, the duodenum, together with its dorsal mesentery and an appreciable part of the pancreas, swings to the right and fuses to the body wall. Secondary fusion of the duodenum to the body wall, massive growth of the liver in the ventral mesentery, and fusion of the superior surface of the liver to the diaphragm restrict the opening to the space enclosed by the ballooned dorsal mesentery associated with the stomach. This restricted opening is the omental foramen, epiploic foramen. The part of the abdominal cavity enclosed by the expanded dorsal mesentery and posterior to the stomach is the omental bursa lesser sac. Access through the omental foramen to this space from the rest of the peritoneal cavity greater sac is inferior to the free edge of the ventral mesentery. Part of the dorsal mesentery that initially forms part of the lesser sac greatly enlarges in an inferior direction, and the two opposing surfaces of the mesentery fuse to form an apron-like structure, the greater omentum. The greater omentum is suspended from the greater curvature of the stomach, lies over other viscera in the abdominal cavity, and is the first structure observed when the abdominal cavity is opened anteriorly. Development of the midgut. The midgut develops into the distal part of the duodenum and the jejunum, ileum, ascending colon, and proximal 2/3 of the transverse colon. A small yolk sac projects anteriorly from the developing midgut into the umbilicus. Rapid growth of the gastrointestinal system results in a loop of the midgut herniating out of the abdominal cavity and into the umbilical cord. As the body grows in size and the connection with the yolk sac is lost, the midgut returns to the abdominal cavity. While this process is occurring, the two limbs of the midgut loop rotate counterclockwise. Figure 4.13, a series A to H, showing the development of the gut mesenteries around their combined central axis, and the part of the loop that becomes the cecum descends into the inferior right aspect of the cavity. The superior mesenteric artery, which supplies the midgut, is at the center of the axis of rotation. The cecum remains intraperitoneal. The ascending colon fuses with the body wall, becoming secondarily retroperitoneal, and the transverse colon remains suspended by its dorsal mesentery, transverse mesocolon. The greater omentum hangs over the transverse colon and the mesocolon and usually fuses with these structures. Development of the hindgut. The distal 1/3 of the transverse colon, descending colon, sigmoid colon, and superior part of the rectum develop from the hindgut. Proximal parts of the hindgut swing to the left and become the descending colon and sigmoid colon. The descending colon and its dorsal mesentery fuse to the body wall, while the sigmoid colon remains intraperitoneal. The sigmoid colon passes through the pelvic inlet and is continuous with the rectum at the level of vertebra C. Skin and muscles of the anterior and lateral abdominal wall and thoracic intercostal nerves. The anterior rami of thoracic spinal nerves, T7 and T12, follow the inferior slope of the lateral parts of the ribs and cross the costal margin to enter the abdominal wall. Figure 4.14. Intercostal nerves T7 to T11 supply skin and muscle of the abdominal wall, as does the subcostal nerve T12. In addition, T5 and T6 supply upper parts of the external oblique muscle of the abdominal wall. T6 also supplies cutaneous innervation to skin over the xiphoid. Skin and muscle in the inguinal and suprapubic regions of the abdominal wall are innervated by L1 and not by thoracic nerves. Figure 4.14, innervation of the anterior abdominal wall. Dermatomes of the anterior abdominal wall are indicated in figure 4.14. In the midline, skin over the infrasternal angle is T6 and that around the umbilicus is T10. L1 innervates skin in the inguinal and suprapubic regions. Muscles of the abdominal wall are innervated segmentally in patterns that generally reflect the patterns of the overlying dermatomes. The groin is a weak area in the anterior abdominal wall. During development, the gonads in both sexes descend from their sites of origin on the posterior abdominal wall into the pelvic cavity in women and the developing scrotum in men, figure 4.15. Before descent, a cord of tissue, the gubernaculum, passes through the anterior abdominal wall and connects the inferior pole of each gonad with primordia of the scrotum in men and the labia majora in women, labioscrotal swellings. A tubular extension, the processus vaginalis, of the peritoneal cavity and the accompanying muscular layers of the anterior abdominal wall project along the gubernaculum on each side into the labioscrotal swellings. In men, the testis, together with its neurovascular structures and its efferent duct, the ductus deferens, descends into the scrotum along a path initially defined by the gubernaculum between the processus vaginalis and the accompanying coverings derived from the abdominal wall. All that remains of the gubernaculum is a connective tissue remnant that attaches the caudal pole of the testis to the scrotum. The inguinal canal is the passage through the anterior abdominal wall created by the processus vaginalis. The spermatic cord is the tubular extension of the layers of the abdominal wall into the scrotum that contains all structures passing between the testis and the abdomen. The distal sac-like terminal end of the spermatic cord on each side contains the testis, associated structures, and the now isolated part of the peritoneal cavity, the cavity of the tunica vaginalis. In women, the gonads descend to a position just inside the pelvic cavity and never pass through the anterior abdominal wall. As a result, the only major structure passing through the inguinal canal is a derivative of the gubernaculum, the round ligament of the uterus. In both men and women, the groin inguinal region is a weak area in the abdominal wall, figure 4.15, and is the site of inguinal hernias, vertebral level Lee. The transpyloric plane is a horizontal plane that transects the body through the lower aspect of vertebra Lee, figure 4.16. It is about midway between the jugular notch and the pubic symphysis and crosses the costal margin on each side at roughly the 9th costal cartilage and crosses through the opening of the stomach into the duodenum, the pyloric orifice, which is just to the right of the body of Lee. The duodenum then makes a characteristic C-shaped loop on the posterior abdominal wall and crosses the midline to open into the jejunum just to the left of the body of vertebra Lee, whereas the head of the pancreas is enclosed by the loop of the duodenum, and the body of the pancreas extends across the midline to the left, and crosses through the body of the pancreas and approximates the position of the hela of the kidneys, though because the left kidney is slightly higher than the right, the transpyloric plane crosses through the inferior aspect of the left hilum and the superior part of the right hilum. The gastrointestinal system and its derivatives are supplied by 3 major arteries. 3 large unpaired arteries branch from the anterior surface of the abdominal aorta to supply the abdominal part of the gastrointestinal tract and all of the structures, liver, pancreas, and gallbladder, to which this part of the gut gives rise during development, figure 4.17. These arteries pass through derivatives of the dorsal and ventral mesenteries to reach the target viscera. These vessels therefore also supply structures such as the spleen and lymph nodes that develop in the mesenteries. These 3 arteries are the celiac artery, which branches from the abdominal aorta at the upper border of vertebra Lee and supplies the foregut, the superior mesenteric artery, which arises from the abdominal aorta at the lower border of vertebra Lee and supplies the midgut, and then the inferior mesenteric artery, which branches from the abdominal aorta at approximately vertebral level LII and supplies the hindgut. Venous shunts from left to right, all blood returning to the heart from regions of the body other than the lungs, flows into the right atrium of the heart. The inferior vena cava is the major systemic vein in the abdomen and drains this region together with the pelvis perineum and both lower limbs, Figure 4.18. The inferior vena cava lies to the right of the vertebral column and penetrates the central tendon of the diaphragm at approximately vertebral level TII. A number of large vessels cross the midline to deliver blood from the left side of the body to the inferior vena cava. One of the most significant is the left renal vein, which drains the kidney, suprarenal gland, and gonad on the same side, abdomen. Another is the left common iliac vein, which crosses the midline at approximately vertebral level LV to join with its partner on the right to form the inferior vena cava. These veins drain the lower limbs, the pelvis, the perineum, and parts of the abdominal wall. And other vessels crossing the midline include the left lumbar veins, which drain the back and posterior abdominal wall on the left side. All venous drainage from the gastrointestinal system passes through the liver. Blood from abdominal parts of the gastrointestinal system and the spleen passes through a second vascular bed in the liver before ultimately returning to the heart. Figure 4.19. Venous blood from the digestive tract, pancreas, gallbladder, and spleen enters the inferior surface of the liver through the large hepatic portal vein. This vein then ramifies like an artery to distribute blood to small endothelial-lined hepatic sinusoids, which form the vascular exchange network of the liver. After passing through the sinusoids, the blood collects in a number of short hepatic veins, which drain into the inferior vena cava just before the inferior vena cava penetrates the diaphragm and enters the right atrium of the heart. Normally, vascular beds drained by the hepatic portal system interconnect through small veins with beds drained by systemic vessels, which ultimately connect directly with either the superior or inferior vena cava. Portocaval anastomosis. Among the clinically most important regions of overlap between the portal and caval systems are those at each end of the abdominal part of the gastrointestinal system, around the inferior end of the esophagus, around the inferior part of the rectum. Small veins that accompany the degenerate umbilical vein round ligament of the liver establish another important portocaval anastomosis. The round ligament of the liver connects the umbilicus of the interior abdominal wall with the left branch of the portal vein as it enters the liver. The small veins that accompany this ligament form a connection between the portal system and para-umbilical regions of the abdominal wall, which drain into systemic veins. Other regions where portal and caval systems interconnect include where the liver is in direct contact with the diaphragm, the bare area of the liver, where the wall of the gastrointestinal tract is in direct contact with the posterior abdominal wall, retroperitoneal areas of the large and small intestine, and the posterior surface of the pancreas. Much of the pancreas is secondarily retroperitoneal. Blockage of the hepatic portal vein or of vascular channels in the liver. Blockage of the hepatic portal vein or of vascular channels in the liver can affect the pattern of venous return from abdominal parts of the gastrointestinal system. Vessels that interconnect the portal and caval systems can become greatly enlarged and tortuous, allowing blood in tributaries of the portal system to bypass the liver, enter the caval system, and thereby return to the heart. Portal hypertension can result in esophageal and rectal varices and in caput medusae, in which systemic vessels that radiate from para-umbilical veins enlarge and become visible on the abdominal wall. Abdominal viscera are supplied by a large prevertebral plexus. Innervation of the abdominal viscera is derived from a large prevertebral plexus associated mainly with the anterior and lateral surfaces of the aorta. Figure 4.20. Branches are distributed to target tissues along vessels that originate from the abdominal aorta. The prevertebral plexus contains sympathetic, parasympathetic, and visceral sensory components, and sympathetic components originate from spinal cord levels T5 to L2. Parasympathetic components are from the vagus nerve X and spinal cord levels S2 to S4. Visceral sensory fibers generally parallel the motor pathways. Regional anatomy. The abdomen is the part of the trunk inferior to the thorax, figure 4.21. Its muscular membranous walls surround a large cavity, the abdominal cavity, which is bounded superiorly by the diaphragm and inferiorly by the pelvic inlet. The abdominal cavity may extend superiorly as high as the fourth intercostal space, and is continuous inferiorly with the pelvic cavity. It contains the peritoneal cavity and the abdominal viscera. Surface topography. Topographical divisions of the abdomen are used to describe the location of abdominal organs and the pain associated with abdominal problems. The two schemes most often used are a 4-quadrant pattern and a 9-region pattern, 4-quadrant pattern. A horizontal transumbilical plane passing through the umbilicus and the intervertebral disc between vertebrae and live, and intersecting with the vertical median plane divides the abdomen into 4 quadrants, the right upper, right lower, and left lower quadrants. Figure 4.22. Figure 4.21 boundaries of the abdominal cavity. Figure 4.22 4-quadrant topographical pattern. 9-region pattern. The 9-region pattern is based on 2 horizontal and 2 vertical planes. Figure 4.23. The superior horizontal plane, the subcostal plane, is immediately inferior to the costal margins, which places it at the lower border of the costal cartilage of rib X and passing posteriorly through the body of vertebra I. Note, however, that sometimes the transpyloric plane, halfway between the jugular notch and the symphysis pubis, or halfway between the umbilicus and the inferior end of the body, of the sternum, passing posteriorly through the lower border of vertebra Li and intersecting with the costal margin at the ends of the 9th costal cartilages, is used instead. The inferior horizontal plane, the intertubercular plane, connects the tubercles of the iliac crests, which access to the abdomen and its contents is usually obtained through incisions in the anterior abdominal wall. Traditionally, incisions have been placed at and around the region of surgical interest. The size of these incisions was usually large to allow good access and optimal visualization of the abdominal cavity. As anesthesia has developed and muscle-relaxing drugs have become widely used, the abdominal incisions have become smaller, are palpable structures 5 centimeters posterior to the anterior superior iliac spines, and passes through the upper part of the body of vertebra LV. The vertical planes pass from the midpoint of the clavicles inferiorly to a point midway between the anterior superior iliac spine and pubic symphysis. These 4 planes establish the topographical divisions in the 9-region organization. The following designations are used for each region: superiorly the right hypochondrium, the epigastric region, and the left hypochondrium; inferiorly the right groin inguinal region, pubic region, and left groin inguinal region; and in the middle the right flank lateral region, the umbilical region, and the left flank lateral region. Figure 4.23. In the clinic, surgical incisions. Currently, the most commonly used large abdominal incision is a central craniocaudate incision from the xiphoid process to the symphysis pubis, which provides wide access to the whole of the abdominal contents and allows an exploratory procedure to be performed, laparotomy. Figure 4.239 region organizational pattern. In the clinic, laparoscopic surgery. Laparoscopic surgery, also known as minimally invasive or keyhole surgery, is performed by operating through a series of small incisions no more than 1 to 2 centimeters in length. As the incisions are much smaller than those used in traditional abdominal surgery, patients experience less postoperative pain and have shorter recovery times. There is also a favorable cosmetic outcome with smaller scars. Several surgical procedures such as appendectomy, cholecystectomy, and hernia repair, as well as numerous orthopedic, urological, and gynecological procedures, are now commonly performed laparoscopically. During the operation, a camera known as a laparoscope is used to transmit live magnified images of the surgical field to a monitor viewed by the surgeon. The camera is inserted into the abdominal cavity through a small incision called a port site, usually at the umbilicus. In order to create enough space to operate, the abdominal wall is elevated by inflating the cavity with gas, typically carbon dioxide. Other long, thin surgical instruments are then introduced through additional port sites, which can be used by the surgeon to operate. The placement of these port sites is carefully planned to allow optimal access to the surgical field. Laparoscopic surgery has been further enhanced with the use of surgical robots. Using these systems, the surgeon moves the surgical instruments indirectly by controlling robotic arms, which are inserted into the operating field through small incisions. Robot-assisted surgery is now routinely used worldwide and has helped overcome some of the limitations of laparoscopy by enhancing the surgeon's dexterity. The robotic system is precise, provides the surgeon with a 3D view of the surgical field, and allows improved degree of rotation and manipulation of the surgical instruments. Several procedures such as prostatectomy and cholecystectomy can now be performed with this method. Laparoscopic single-site surgery, also known as single-port laparoscopy, is the most recent advance in laparoscopic surgery. This method uses a single incision, usually umbilical, to introduce a port with several operating channels and can be performed with or without robotic assistance. Benefits include less postoperative pain, a faster recovery time, and an even better cosmetic result than traditional laparoscopic surgery. Abdominal wall. The abdominal wall covers a large area. It is bounded superiorly by the xiphoid process and costal margins, posteriorly by the vertebral column, and inferiorly by the upper parts of the pelvic bones. Its layers consist of skin, superficial fascia, subcutaneous tissue, muscles and their associated deep fascias, extraperitoneal fascia, and parietal perineum, figure 4.24. Superficial fascia. The superficial fascia of the abdominal wall, subcutaneous tissue of abdomen, is a layer of fatty connective tissue. It is usually a single layer similar to and continuous with the superficial fascia throughout other regions of the body. However, in the lower region of the anterior part of the abdominal wall, below the umbilicus, it forms two layers, a superficial fatty layer and a deeper membranous layer, superficial layer. The superficial fatty layer of superficial fascia, Camper's fascia, contains fat and varies in thickness, figs 4.25 and 4.26. It is continuous over the inguinal ligament with the superficial fascia of the thigh and with a similar layer in the perineum. In men, this superficial layer continues over the penis and, after losing its fat and fusing with the deeper layer of superficial fascia, continues into the scrotum, where it forms a specialized fascial layer containing smooth muscle fibers, the dartos fascia. In women, this superficial layer retains some fat and is a component of the labia majora, deeper layer. The deeper membranous layer of superficial fascia, scarpa's fascia, is thin and membranous and contains little or no fat, figure 4.25. Inferiorly, it continues into the thigh, but just below the inguinal ligament, it fuses with the deep fascia of the thigh, the fascia lata, figure 4.26. In the midline, it is firmly attached to the linea alba and the symphysis pubis. It continues into the anterior part of the perineum, where it is firmly attached to the ischiopubic rami and to the posterior margin of the perineal membrane. Here it is referred to as the superficial perineal fascia, Cole's fascia. In men, the deeper membranous layer of superficial fascia blends with the superficial layer as they both pass over the penis, forming the superficial fascia of the penis before they continue into the scrotum, where they form the dartos fascia, figure 4.25. Also, in men, extensions of the deeper membranous layer of superficial fascia attached to the pubic symphysis pass inferiorly onto the dorsum and sides of the penis to form the fundiform ligament of penis. In women, The membranous layer of the superficial fascia continues into the labia majora and the anterior part of the perineum. Anterolateral muscles. There are 5 muscles in the anterolateral group of abdominal wall muscles. 3 flap muscles whose fibers begin posterolaterally, pass anteriorly, and are replaced by an aponeurosis as the muscle continues toward the midline. The external oblique, internal oblique, and transversus abdominis muscles. 2 vertical muscles near the midline, which are enclosed within a tendinous sheath formed by the aponeuroses of the flap muscles, the rectus abdominis and pyramidalis muscles. Each of these 5 muscles has specific actions, but together the muscles are critical for the maintenance of many normal physiological functions. By their positioning, they form a firm but flexible wall that keeps the abdominal viscera within the abdominal cavity, protects the viscera from injury, and helps maintain the position of the viscera in the erect posture against the action of gravity. In addition, contraction of these muscles assists in both quiet and forced expiration by pushing the viscera upward, which helps push the relaxed diaphragm further into the thoracic cavity, and in coughing and vomiting. All these muscles are also involved in any action that increases intra-abdominal pressure, including parturition, childbirth, micturition urination, and defecation expulsion of feces from the rectum. Flap muscles, external oblique. The most superficial of the 3 flap muscles in the anterolateral group of abdominal wall muscles is the external oblique, which is immediately deep to the superficial fascia. Figure 4.27, Table 4.1. Its laterally placed muscle fibers pass in an inferomedial direction, while its large, aponeurotic component covers the anterior part of the abdominal wall to the midline. Approaching the midline, the aponeuroses are entwined, forming the linea alba, which extends from the xiphoid process to the pubic symphysis. Associated ligaments. The lower border of the external oblique, aponeurosis, forms the inguinal ligament on each side. Figure 4.27. This thickened, reinforced free edge of the external oblique aponeurosis passes between the anterior superior iliac spine laterally and the pubic tubercle medially. Figure 4.28. It folds under itself, forming a trough, which plays an important role in the formation of the inguinal canal. Several other ligaments are also formed from extensions of the fibers at the medial end of the inguinal ligament. The lacunar ligament is a crescent-shaped extension of fibers at the medial end of the inguinal ligament that pass backward to attach to the pecten pubis on the superior ramus of the pubic bone. Figs 4.28 and 4.29. Figure 4.2. 8 ligaments formed from the external oblique aponeurosis. Additional fibers extend from the lacunar ligament along the pecten pubis of the pelvic brim to form the pectineal Cooper's ligament. Internal oblique. Deep to the external oblique muscle is the internal oblique muscle, which is the second of the 3 flap muscles. Figure 4.30, Table 4.1. This muscle is smaller and thinner than the external oblique, with most of its muscle fibers passing in a superomedial direction. Its lateral muscular components end anteriorly as an aponeurosis that blends into the linea alba at the midline. Transversus abdominis. Deep to the internal oblique muscle is the transversus abdominis muscle. Figure 4.31, Table 4.1, so named because of the direction of most of its muscle fibers. It ends in an anterior aponeurosis, which blends with the linea alba at the midline. Fig. Transversalis fascia. Each of the 3 flat muscles is covered on its anterior and posterior surfaces by a layer of deep or investing fascia. In general, these layers are unremarkable, except for the layer deep to the transversus abdominis muscle, the transversalis fascia, which is better developed. The transversalis fascia is a continuous layer of deep fascia that lines the abdominal cavity and continues into the pelvic cavity. It crosses the midline anteriorly, associating with the transversalis fascia of the opposite side, and is continuous with the fascia on the inferior surface of the diaphragm. It is continuous posteriorly with the deep fascia, covering the muscles of the posterior abdominal wall and attaches to the thoracolumbar fascia. After attaching to the crest of the ilium, the transversalis fascia blends with the fascia covering the muscles associated with the upper regions of the pelvic bones and with similar fascia covering the muscles of the pelvic cavity. At this point, it is referred to as the parietal pelvic or endopelvic fascia. There is therefore a continuous layer of deep fascia surrounding the abdominal cavity that is thick in some areas, thin in others, attached or free, and participates in the formation of specialized structures. Vertical muscles. Rectus abdominis. The two vertical muscles in the anterolateral group of abdominal wall muscles are the large rectus abdominis and the small pyramidalis, figure 4.3.2, table 4.1. The rectus abdominis is a long, flat muscle and extends the length of the anterior abdominal wall. It is a paired muscle, separated in the midline by the linea alba, and it, table 4.1, abdominal wall muscles. Muscle external oblique, internal oblique transversus abdominis, rectus abdominis pyramidalis origin. Muscular slips from the outer surfaces of the lower 8 ribs, ribs V to chi and thoracolumbar fascia. Iliac crest between origins of external and transversus. Lateral 2/3 of inguinal ligament thoracolumbar fascia. Medial lip of iliac crest. Lateral 1/3 of inguinal ligament. Costal cartilages lower. 6 ribs, ribs 7 to chi. Pubic crest, pubic tubercle, and pubic symphysis front of pubis and pubic symphysis insertion, lateral lip of iliac crest, aponeurosis ending in midline raphe linea alba, inferior border of the lower 3 or 4 ribs, aponeurosis ending in linea alba, pubic crest and pectineal line aponeurosis ending in linea alba, pubic crest and pectineal line costal cartilages of ribs V to 7. Xiphoid process into linea alba innervation anterior rami of lower 6 thoracic spinal nerves. T7 to T12 anterior rami of lower 6 thoracic spinal nerves. T7 to T12 and L1 anterior rami of lower 6 thoracic spinal nerves. T7 to T12 and L1 anterior rami of lower 7 thoracic spinal nerves. T7 to T12 anterior ramus of T12 function, compress abdominal contents, both muscles flex trunk, each muscle bends trunk to same side, turning anterior part of abdomen to opposite side, compress abdominal contents, both muscles flex trunk, each muscle bends trunk and turns anterior part of abdomen to same side, compress abdominal contents, flex vertebral column, tense abdominal wall tenses the linea alba, widens and thins as it ascends from the pubic symphysis to the costal margin. Along its course, it is intersected by 3 or 4 transverse fibrous bands or tendinous intersections, figure 4.32. These are easily visible on individuals with well-developed rectus abdominis muscles, pyramidalis. The second vertical muscle is the pyramidalis. This small triangular muscle, which may be absent, is anterior to the rectus abdominis and has its base on the pubis, and its apex is attached superiorly and medially to the linea alba, figure 4.32, rectus sheath. The rectus abdominis and pyramidalis muscles are enclosed in an aponeurotic tendinous sheath, the rectus sheath formed by a unique layering of the aponeuroses of the external and internal oblique and transversus abdominis muscles, figure 4.33. The rectus sheath completely encloses the upper 3/4 of the rectus abdominis and covers the anterior surface of the lower 1/4 of the muscle. As no sheath covers the posterior surface of the lower quarter of the rectus abdominis muscle, the muscle at this point is in direct contact with the transversalis fascia. The formation of the rectus sheath surrounding the upper 3/4 of the rectus abdominis muscle has the following pattern. The anterior wall consists of the aponeurosis of the external oblique and half of the aponeurosis of the internal oblique, which splits at the lateral margin of the rectus abdominis. The posterior wall of the rectus sheath consists of the other half of the aponeurosis of the internal oblique and the aponeurosis of the transversus abdominis. At a point midway between the umbilicus and the pubic symphysis, corresponding to the beginning of the lower 1/4 of the rectus abdominis muscle, all of the aponeuroses move anterior to the rectus muscle. There is no posterior wall of the rectus sheath, and the anterior wall of the sheath consists of the aponeuroses of the external oblique, the internal oblique, and the transversus abdominis muscles. From this point inferiorly, the rectus abdominis muscle is in direct contact with the transversalis fascia. Marking this point of transition is an arch of fibers. The arcuate line, see Figure 4.32, Figure 4.3, reorganization of the rectus sheath. A, transverse section through the upper 3/4 of the rectus sheath. B, transverse section through the lower 1/4 of the rectus sheath. Extraperitoneal fascia. Deep to the transversalis fascia is a layer of connective tissue, the extraperitoneal fascia, which separates the transversalis fascia from the peritoneum, Figure 4.34. Containing varying amounts of fat, this layer not only lines the abdominal cavity, but is also continuous with a similar layer lining the pelvic cavity. It is abundant on the posterior abdominal wall, especially around the kidneys, continues over organs covered by peritoneal reflections, and, as the vasculature is located in this layer, extends into mesenteries with the blood vessels. Viscera in the extraperitoneal fascia are referred to as retroperitoneal. In the description of specific surgical procedures, the terminology used to describe the extraperitoneal fascia is further modified. The fascia toward the anterior side of the body is described as preperitoneal, or less commonly, properitoneal, and the fascia toward the posterior side of the body has been described as retroperitoneal, Figure 4.35. Examples of the use of these terms would be the continuity of fat in the inguinal canal with the preperitoneal fat and a transabdominal preperitoneal laparoscopic repair of an inguinal hernia, peritoneum. Deep to the extraperitoneal fascia is the peritoneum, see Figs 4.6 and 4.7 on pp. 260 to 261. This thin serous membrane lines the walls of the abdominal cavity and at various points reflects onto the abdominal viscera, providing either a complete or a partial covering. The peritoneum lining the walls is the parietal peritoneum. The peritoneum covering the viscera is the visceral peritoneum. The continuous lining of the abdominal walls by the parietal peritoneum forms a sac. This sac is closed in men but has 2 openings in women where the uterine tubes provide a passage to the outside. The closed sac in men and the semi-closed sac in women is called the peritoneal cavity. 284, Figure 4.34 transverse section, showing the layers of the abdominal wall. Innervation. The skin, muscles, and parietal peritoneum of the anterolateral abdominal wall are supplied by T7 to T12 and L1 spinal nerves. The anterior rami of these spinal nerves pass around the body from posterior to anterior in an inframedial direction, Figure 4.36. As they proceed, they give off a lateral cutaneous branch and end as an anterior cutaneous branch. The intercostal nerves, 7 to T11, leave their intercostal spaces, passing deep to the costal cartilages, continue onto the anterolateral abdominal wall between the internal oblique and transversus abdominis muscles, Figure 4.37. Reaching the lateral edge of the rectus sheath, they enter the rectus sheath and pass posterior to the lateral aspect of the rectus abdominis muscle. Approaching the midline, an anterior cutaneous branch passes through the rectus abdominis muscle and the anterior wall of the rectus sheath to supply the skin. Figure 4.36. Innervation of the anterolateral abdominal wall. Figure 4.37. Path taken by the nerves innervating the anterolateral abdominal wall. Spinal nerve. T12. The subcostal nerve follows a similar course as the intercostals. Branches of L1, the iliohypogastric nerve and ilioinguinal nerve, which originate from the lumbar plexus, follow similar courses initially, but deviate from this pattern near their final destination. Along their course, nerves T7 to T12 and L1 supply branches to the anterolateral abdominal wall muscles and the underlying parietal peritoneum. All terminate by supplying skin, and nerves T7 to T9 supply the skin from the xiphoid process to just above the umbilicus. Indeed, T10 supplies the skin around the umbilicus. T11, T12, and L1 supply the skin from just below the umbilicus to and including the pubic region, figure 4.38. Additionally, the ilioinguinal nerve, a branch of L1, supplies the anterior surface of the scrotum or labia majora and sends a small cutaneous branch to the thigh. Figure 4.38 dermatomes of the anterolateral abdominal wall. Arterial supply and venous drainage. Numerous blood vessels supply the anterolateral abdominal wall superficially. On the superior part of the wall is supplied by branches from the musculophrenic artery, a terminal branch of the internal thoracic artery, and the inferior part of the wall is supplied by the medially placed superficial epigastric artery and the laterally placed superficial circumflex iliac artery, both branches of the femoral artery, figure 4.39. At a deeper level, the superior part of the wall is supplied by the superior epigastric artery, a terminal branch of the internal thoracic artery, and the lateral part of the wall is supplied by branches of the 10th and 11th intercostal arteries and the subcostal artery, and the inferior part of the wall is supplied by the medially placed inferior epigastric artery and the laterally placed deep circumflex iliac artery, both branches of the external iliac artery, figure 4.39, arterial supply to the anterolateral abdominal wall. The superior and inferior epigastric arteries both enter the rectus sheath. They are posterior to the rectus abdominis muscle throughout their course, and anastomose with each other, figure 4.40. Veins of similar names follow the arteries and are responsible for venous drainage. Lymphatic drainage. Lymphatic drainage of the anerolateral abdominal wall follows the basic principles of lymphatic drainage. Superficial lymphatics above the umbilicus pass in a superior direction to the axillary nodes, while drainage below the umbilicus passes in an inferior direction to the superficial inguinal nodes. Deep lymphatic drainage follows the deep arteries back to peristernal nodes along the internal thoracic artery, lumbar nodes along the abdominal aorta, and external iliac nodes along the external iliac artery. Groin. The groin inguinal region is the area of junction between the anterior abdominal wall and the thigh. In this area, the abdominal wall is weakened from changes that occurred during development, and a peritoneal sac or diverticulum, with or without abdominal contents, can therefore protrude through it, creating an inguinal hernia. This type of hernia can occur in both sexes, but it is most common in males. The inherent weakness in the anterior abdominal wall and the groin is caused by changes that occurred during the development of the gonads. Before the descent of the testes and ovaries from their initial position high in the posterior abdominal wall, a peritoneal outpouching, the processus vaginalis, forms, figure 4.41, protruding through the various layers of the interior abdominal wall and acquiring coverings from each. The transversalis fascia forms its deepest covering. The second covering is formed by the musculature of the internal oblique. A covering from the transversus abdominis muscle is not acquired because the processus vaginalis passes under the arching fibers of this abdominal wall muscle. Its most superficial covering is the aponeurosis of the external oblique. As a result, the processus vaginalis is transformed into a tubular structure with multiple coverings from the layers of the anterior abdominal wall. This forms the basic structure of the inguinal canal. The final event in this development is the descent of the testes into the scrotum or of the ovaries into the pelvic cavity. This process depends on the development of the gubernaculum, which extends from the inferior border of the developing gonad to the labioscrotal swellings, figure 4.41. The processus vaginalis is immediately anterior to the gubernaculum within the inguinal canal. In men, as the testes descend, the testes and their accompanying vessels, ducts, and nerves pass through the inguinal canal, and are therefore surrounded by the same fascial layers of the abdominal wall. Testicular descent completes the formation of the spermatic cord in men. Figure 4.4. One descent of the testis from week 7 post-fertilization to birth. In women, the ovaries descend into the pelvic cavity and become associated with the developing uterus. Therefore, the only remaining structure passing through the inguinal canal is the round ligament of the uterus, which is a remnant of the gubernaculum. The development sequence is concluded in both sexes when the processus vaginalis obliterates. If this does not occur or is incomplete, a potential weakness exists in the anterior abdominal wall, and an inguinal hernia may develop. In males, only proximal regions of the processus vaginalis obliterate. The distal end expands to enclose most of the testis in the scrotum. In other words, the cavity of the tunica vaginalis in men forms as an extension of the developing peritoneal cavity that becomes separated off during development. Inguinal canal. The inguinal canal is a slit-like passage that extends in a downward and medial direction just above and parallel to the lower half of the inguinal ligament. It begins at the deep inguinal ring and continues for approximately 4 centimeters, ending at the superficial inguinal ring, figure 4.42. The contents of the canal are the genital branch of the genitofemoral nerve, the spermatic cord in men, and the round ligament of the uterus in women. Additionally, in both sexes, the ilioinguinal nerve passes through part of the canal, exiting through the superficial inguinal ring with the other contents. Deep inguinal ring. The deep internal inguinal ring is the beginning of the inguinal canal and is at a point midway between the anterior superior iliac spine and the pubic symphysis, figure 4.43. It is just above the inguinal ligament and immediately lateral to the inferior epigastric vessels, although sometimes referred to as a defect or opening in the transversalis fascia. It is actually the beginning of the tubular evagination of transversalis fascia that forms one of the coverings, the internal spermatic fascia of the spermatic cord in men, or the round ligament of the uterus in women. Superficial inguinal ring. The superficial external inguinal ring is the end of the inguinal canal and is superior to the pubic tubercle, figure 4.44. It is a triangular opening in the aponeurosis of the external oblique, with its apex pointing superolaterally and its base formed by the pubic crest. The 2 remaining sides of the triangle, the medial crus and the lateral crus, are attached to the pubic symphysis and a pubic tubercle respectively. At the apex of the triangle, the 2 crura are held together by crossing intercrural fibers, which prevent further widening of the superficial ring. As with the deep inguinal ring, the superficial inguinal ring is actually the beginning of the tubular evagination of the aponeurosis of the external oblique onto the structures traversing the inguinal canal and emerging from the superficial inguinal ring. This continuation of tissue over the spermatic cord is the external spermatic fascia. Figure 4.44 superficial inguinal ring and the aponeurosis of the external oblique. Abdomen. Anterior wall. The anterior wall of the inguinal canal is formed along its entire length by the aponeurosis of the external oblique muscle, figure 4.44. It is also reinforced laterally by the lower fibers of the internal oblique that originate from the lateral 2/3 of the inguinal ligament, figure 4.5. This adds an additional covering over the deep inguinal ring, which is a potential point of weakness in the anterior abdominal wall. Furthermore, as the internal oblique muscle covers the deep inguinal ring, it also contributes a layer, the cremasteric fasciae containing the cremasteric muscle, to the coverings of the structures traversing the inguinal canal. Posterior wall. The posterior wall of the inguinal canal is formed along its entire length by the transversalis fascia See Figure 4.43. It is reinforced along its medial 1/3 by the conjoint tendon inguinal falx, Figure 4.45. This tendon is the combined insertion of the transversus abdominis and internal oblique muscles into the pubic crest and pectineal line. As with the internal oblique muscles reinforcement of the area of the deep inguinal ring, the position of the conjoint tendon posterior to the superficial inguinal ring provides additional support to a potential point of weakness in the anterior abdominal wall, roof. The roof superior wall of the inguinal canal is formed by the arching fibers of the transversus abdominis and internal oblique muscles figs 4.45 and 4.46. They pass from their lateral points of origin from the inguinal ligament to their common medial attachment as the conjoint tendon. Floor. The floor inferior wall of the inguinal canal is formed by the medial 1/2 of the inguinal ligament. This rolled under free margin of the lowest part of the aponeurosis of the external oblique forms a gutter or trough on which the contents of the inguinal canal are positioned. The lacunar ligament reinforces most of the medial part of the gutter. Contents. The contents of the inguinal canal are the spermatic cord in men and the round ligament of the uterus and genital branch of the genitofemoral nerve in women. Figure 4.4, 6 transversus abdominis muscle and the inguinal canal. These structures enter the inguinal canal through the deep inguinal ring and exit through the superficial inguinal ring. Additionally, the ilioinguinal nerve L1 passes through part of the inguinal canal. This nerve is a branch of the lumbar plexus, enters the abdominal wall posteriorly by piercing the internal surface of the transversus abdominis muscle, and continues through the layers of the anterior abdominal wall by piercing the internal oblique muscle. As it continues to pass inframedially, it enters the inguinal canal. It continues down the canal to exit through the superficial inguinal ring. Spermatic cord. The spermatic cord begins to form proximally at the deep inguinal ring and consists of structures passing between the abdominopelvic cavities and the testis and the 3 fascial coverings that enclose these structures. Figure 4.47. The structures in the spermatic cord include the ductus deferens, the testicular to the ductus deferens from the inferior vesical artery, the testicular artery from the abdominal aorta, the pampiniform plexus of veins, testicular veins, pronatend, the cremasteric artery and vein, small vessels associated with the cremasteric fascia, the genital branch of the genitofemoral nerve, innervation to the cremasteric muscle, sympathetic and visceral afferent nerve fibers, emphatics, and remnants of the processus vaginalis. These structures enter the deep inguinal ring, proceed down the inguinal canal, and exit from the superficial inguinal ring, having acquired the 3 fascial coverings during their journey. This collection of structures and fascias continues into the scrotum, where the structures connect with the testes and the fascias surround the testes. 3 fascias enclose the contents of the spermatic cord. Once the internal spermatic fascia, which is the deepest layer, arises from the transversalis fascia and is attached to the margins of the deep inguinal ring. The cremasteric fascia with the associated cremasteric muscle, which is the middle fascial layer, arises from the internal oblique muscle. The external spermatic fascia, which is the most superficial covering of the spermatic cord, arises from the aponeurosis of the external oblique muscle and is attached to the margins of the superficial inguinal ring. Figure 4.47a, round ligament of the uterus. The round ligament of the uterus is a cord-like structure that passes from the uterus to the deep inguinal ring, where it enters the inguinal canal. Figure 4.47b. It passes down the inguinal canal and exits through the superficial inguinal ring. At this point, it is changed from a cord-like structure to a few strands of tissue, which attach to the connective tissue associated with the labia majora. As it traverses the inguinal canal, it acquires the same coverings as the spermatic cord in men. As the round ligament exits the superficial inguinal ring, the coverings are indistinguishable from the tissue strands of the ligament itself. The round ligament of the uterus is the long distal part of the original gubernaculum in the fetus that extends from the ovary to the labioscrotal swellings. From its attachment to the uterus, the round ligament of the uterus continues to the ovary, as the ligament of the ovary that develops from the short proximal end of the gubernaculum, figure 4.47a spermatic cord men. In the clinic, cremasteric reflex. In men, the cremaster muscle and cremasteric fascia form the middle or second covering of the spermatic cord. This muscle and its associated fascia are supplied by the genital branch of the genitofemoral nerve L1-O2. Contraction of this muscle and the resulting elevation of the testis can be stimulated by a reflex arc, gently touching the skin at and around the anterior aspect of the superior part of the thigh, stimulates the sensory fibers in the ilioinguinal nerve. These sensory fibers enter the spinal cord at level L1. At this level, the sensory fibers stimulate the motor fibers carried in the genital branch of the genitofemoral nerve, which results in contraction of the cremaster muscle and elevation of the testis. The cremasteric reflex is more active in children, tending to diminish with age. As with many reflexes, it may be absent in certain neurological disorders. Although it can be used for testing spinal cord function at level L1 in men, its clinical use is limited. Inguinal hernias. An inguinal hernia is the protrusion or passage of a peritoneal sac, with or without abdominal contents, through a weakened part of the abdominal wall in the groin. It occurs because the peritoneal sac enters the inguinal canal either indirectly through the deep inguinal ring or indirectly through the posterior wall of the inguinal canal. Inguinal hernias are therefore classified as either indirect or direct. Indirect inguinal hernias. The indirect inguinal hernia is the most common of the two types of inguinal hernia and is much more common in men than in women, figure 4.48. It occurs because some, part, or all of the embryonic processus vaginalis remains open or patent. It is therefore referred to as being congenital in origin. The protruding peritoneal sac enters the inguinal canal by passing through the deep inguinal ring, just lateral to the inferior epigastric vessels. The extent of its excursion down the inguinal canal depends on the amount of processus vaginalis that remains patent. If the entire processus vaginalis remains patent, the peritoneal sac may traverse the length of the canal, exit the superficial inguinal ring, and continue into the scrotum in men or the labia majus in women. In this case, the protruding peritoneal sac acquires the same three coverings as those associated with the spermatic cord in men or the round ligament of the uterus in women. Direct inguinal hernias. A peritoneal sac that enters the medial end of the inguinal canal directly through a weakened posterior wall is a direct inguinal hernia, figure 4.49. It is usually described as acquired because it develops when abdominal musculature has been weakened and is commonly seen in mature men. The bulging occurs medial to the inferior epigastric vessels in the inguinal triangle, Hesselbach's triangle, which is bounded laterally by the inferior epigastric artery, medially by the rectus abdominis muscle, and inferiorly by the inguinal ligament, figure 4.50. Internally, a thickening of the transversalis fascia, the iliopubic tract, follows the course of the inguinal ligament, figure 4.50. A direct inguinal hernia does not traverse the entire length of the inguinal canal, but may exit through the superficial inguinal ring. When this occurs, the peritoneal sac acquires a layer of external spermatic fascia and can extend like an indirect hernia into the scrotum. Figure 4.50, Comte laparoscopic view showing the parietal peritoneum still covering the area. In the clinic, masses around the groin Around the groin there is a complex confluence of anatomical structures. Careful examination and good anatomical knowledge allow determination of the correct anatomical structure from which the mass arises, and therefore the diagnosis. The most common masses in the groin are hernias. The key to groin examination is determining the position of the inguinal ligament. The inguinal ligament passes between the anterior superior iliac spine laterally and the pubic tubercle medially. Inguinal hernias are above the inguinal ligament and are usually more apparent on standing. A visual assessment of the lump is necessary, bearing in mind the anatomical landmarks of the inguinal ligament. In men, it is wise to examine the scrotum to check for a lump. If an abnormal mass is present, an inability to feel its upper edge suggests that it may originate from the inguinal canal and might be a hernia. By placing the hand over the lump and asking the patient to cough, the lump bulges outward. An attempt should be made to reduce the swelling by applying gentle, firm pressure over the lump. If the lump is reducible, the hand should be withdrawn, and careful observation will reveal recurrence of the mass. The position of an abnormal mass in the groin relative to the pubic tubercle is very important, as are the presence of increased temperature and pain, which may represent early signs of strangulation or infection. As a general rule, an inguinal hernia appears through the superficial inguinal ring above the pubic tubercle and crest. A femoral hernia, see below, appears through the femoral canal below and lateral to the pubic tubercle. A hernia is the protrusion of a viscus, in part or in whole, through a normal or abnormal opening. The viscus usually carries a covering of parietal peritoneum, which forms the lining of the hernial sac. Inguinal hernias. Hernias occur in a variety of regions. The commonest site is the groin of the lower anterior abdominal wall. In some patients, inguinal hernias are present from birth, congenital, and are caused by the persistence of the processus vaginalis and the passage of viscera through the inguinal canal. Acquired hernias occur in older patients, and causes include raised intra-abdominal pressure, e.g., from repeated coughing associated with lung disease, damage to nerves of the anterior abdominal wall, e.g., from surgical abdominal incisions, and weakening of the walls of the inguinal canal. One of the potential problems with hernias is that bowel and fat may become stuck within the hernial sac. This can cause appreciable pain and bowel obstruction, necessitating urgent surgery. Another potential risk is strangulation of the hernia, in which the blood supply to the bowel is cut off at the neck of the hernial sac, rendering the bowel ischemic and susceptible to perforation. Figure 4. The hernial sac of an indirect inguinal hernia enters the deep inguinal ring and passes through the inguinal canal. If the hernia is large enough, the hernial sac may emerge through the superficial inguinal ring. In men, such a hernia may extend into the scrotum. Figure 4.52. The hernial sac of a direct inguinal hernia pushes forward through the posterior wall of the inguinal canal immediately. In the clinic, Kant. Figure 4.51, coronal CT shows a large inguinal hernia containing loops of large and small bowel arrow on the left side of a male patient, posterior to the superficial inguinal ring. The hernia protrudes directly forward medial to the inferior epigastric vessels and through the superficial inguinal ring. The differentiation between an indirect and a direct inguinal hernia is made during surgery when the inferior epigastric vessels are identified at the medial edge of the deep internal ring. An indirect hernial sac passes lateral to the inferior epigastric vessels. A direct hernia is medial to the inferior epigastric vessels. Inguinal hernias occur more commonly in men than in women, possibly because men have a much larger inguinal canal than women. Figure 4.52 right, indirect inguinal hernia, T2, fat-saturated, weighted magnetic resonance image in the coronal plane of a male groin. Femoral hernias. A femoral hernia passes through the femoral canal and into the medial aspect of the anterior thigh. The femoral canal lies at the medial edge of the femoral sheath, which contains the femoral artery, femoral vein, and lymphatics. The neck of the femoral canal is extremely narrow and is prone to trapping bowel within the SAC, so making this type of hernia irreducible and susceptible to bowel strangulation. Femoral hernias are usually acquired, are not congenital, and most commonly occur in middle-aged and elderly populations. In addition, because women generally have wider pelvises than men, they tend to occur more commonly in women. Sportsman's groin, sportsman's hernia. The groin can loosely be defined as the area where the leg meets the trunk near the midline. Here, the abdominal muscles of the trunk blend in with adductor muscles of the thigh. The medial end of the inguinal ligament attaches to the pubic tubercle. The pubic symphysis attaches the two pubic bones together, and the superficial external inguinal ring occurs. It also is in and around this region where there is considerable translation of force during most athletic and sporting activities. Pain in the groin or pubic region can be due to numerous causes, which include inflammatory changes at the pubic symphysis, insertional problems of the rectus abdominis, adductor longus, and hernias. Continues. In the clinic, Kant. Umbilical hernias. Umbilical hernias are rare. Occasionally they are congenital and result from failure of the small bowel to return to the abdominal cavity from the umbilical cord during development. After birth, umbilical hernias may result from incomplete closure of the umbilicus navel. Overall, most of these hernias close in the first year of life, and surgical repair is not generally attempted until later. Para-umbilical hernias may occur in adults at and around the umbilicus and often have small necks, so requiring surgical treatment. Incisional hernias occur through a defect in the scar of a previous abdominal operation. Usually, the necks of these abdominal viscera, peritoneum, a thin membrane, the peritoneum, lines the walls of the abdominal cavity and covers much of the viscera. The parietal peritoneum lines the walls of the cavity, and the visceral peritoneum covers the viscera. Between the parietal and visceral layers of peritoneum is a potential space, the peritoneal cavity. Abdominal viscera either are suspended in the peritoneal cavity by folds of peritoneum mesenteries or are outside the peritoneal cavity. Organs suspended in the cavity are referred to as intraperitoneal, figure 4.53. Organs outside the peritoneal cavity with only one surface or part of one surface covered by peritoneum are retroperitoneal, innervation of the peritoneum. The parietal peritoneum associated with the abdominal wall is innervated by somatic afferents carried in branches of the associated spinal nerves and is therefore sensitive to well-localized pain. The visceral peritoneum is innervated by visceral afferents that accompany autonomic nerves, sympathetic and parasympathetic, back to the central nervous system. Activation of these fibers can lead to referred and poorly localized sensations of discomfort and to reflex visceral motor activity. Hernias are wide and do not therefore strangulate the viscera they contain. Other hernias. A Spigelian hernia passes upward through the arcuate line into the lateral border at the lower part of the posterior rectus sheath. It may appear as a tender mass on one side of the lower anterior abdominal wall. Abdominopelvic cavity hernias can also develop in association with the pelvic walls, and sites include the obturator canal, the greater sciatic foramen, and above and below the piriformis muscle. Peritoneal cavity. The peritoneal cavity is subdivided into the greater sac and the omental bursa. Lesser sac, figure 4.54. The greater sac accounts for most of the space in the peritoneal cavity, beginning superiorly at the diaphragm and continuing inferiorly into the pelvic cavity. It is entered once the parietal peritoneum has been penetrated. The omental bursa is a smaller subdivision of the peritoneal cavity posterior to the stomach and liver and is continuous with the greater sac through an opening, the omental epiploic foramen, figure 4.55. Surrounding the omental epiploic foramen are numerous structures covered with peritoneum. They include the portal vein, hepatic artery proper, and bile duct anteriorly. the inferior vena cava posteriorly, the caudate lobe of the liver superiorly, and the first part of the duodenum inferiorly, diaphragm, liver, lesser omentum, stomach transverse mesocolon, transverse colon, greater sac, omental bursa pancreas, duodenum, mesentery, greater omentum, small intestine, figure 4.5. 4 greater and lesser sacs of the peritoneal cavity, figure 4.5, transverse section illustrating the continuity between the greater and lesser sacs through the omental epiploic foramen. In the clinic, peritoneum. A small volume of peritoneal fluid within the peritoneal cavity lubricates movement of the viscera suspended in the abdominal cavity. It is not detectable on any available imaging such as ultrasound or computed tomography. In various pathological conditions, e.g. in liver cirrhosis, acute pancreatitis, or heart failure, the volume of peritoneal fluid can increase. This is known as ascites. In cases of high volume of free intraperitoneal fluid, marked abdominal distension can be observed, figure 4.56. The peritoneal space has a large surface area, which facilitates the spread of disease through the peritoneal cavity and over the bowel and visceral surfaces. Conversely, this large surface area can be used for administering certain types of treatment and a number of procedures. Ventriculoperitoneal shunts, patients with obstructive hydrocephalus and excessive accumulation of cerebrospinal fluid within the cerebroventricular system require continuous drainage of this fluid. This is achieved by placing a fine bore catheter through the skull into the cerebral ventricles and placing the extracranial part of the tube beneath the scalp and skin of the neck and chest wall, and then through the abdominal wall into the peritoneal cavity. Cerebrospinal fluid drains through the tube into the peritoneal cavity where it is absorbed. Dialysis and peritoneal dialysis. People who develop renal failure require dialysis to live. There are 2 methods. In the first method, hemodialysis, blood is taken from the circulation, dialyzed through a complex artificial membrane, and returned to the body. A high rate of blood flow is required to remove excess body fluid, exchange electrolytes, and remove noxious metabolites. To accomplish this, either an arteriovenous fistula is established surgically by connecting an artery to a vein, usually in the upper limb, and requiring approximately 6 weeks to mature, and is cannulated each time the patient returns for dialysis, or a large bore cannula is placed into the right atrium through which blood can be aspirated and returned. In the second method, peritoneal dialysis, the peritoneum is used as the dialysis membrane. The large surface area of the peritoneal cavity is an ideal dialysis. Figure 4.56 coronal CT shows ascites fluid in abdominal cavity. Membrane for fluid and electrolyte exchange. To accomplish dialysis, a small tube is inserted through the abdominal wall and dialysis fluid is injected into the peritoneal cavity. Electrolytes and molecules are exchanged across the peritoneum between the fluid and blood. Once dialysis is completed, the fluid is drained. Peritoneal spread of disease. The large surface area of the peritoneal cavity allows infection and malignant disease to spread easily throughout the abdomen. Figure 4.57. If malignant cells enter the peritoneal cavity by direct invasion, e.g. from colon or ovarian cancer, spread may be rapid. Similarly, a surgeon excising a malignant tumor and releasing malignant cells into the peritoneal cavity may cause an appreciable worsening of the patient's prognosis. Infection can also spread across the large surface area. The peritoneal cavity can also act as a barrier to and container of disease. Intra-abdominal infection therefore tends to remain below the diaphragm rather than spread into other body cavities. Perforated bowel. A perforated bowel, e.g. caused by a perforated duodenal ulcer, often leads to the release of gas into the peritoneal cavity. This peritoneal gas can be easily visualized on an erect chest radiograph. Gas can be demonstrated in extremely small amounts beneath the diaphragm. A patient with severe abdominal pain and subdiaphragmatic gas needs a laparotomy, figure 4.58. Figure 4.57 peritoneal metastasis on the surface of the liver. Computed tomogram in the axial plane of the upper abdomen. Figure 4.58 radiograph of subdiaphragmatic gas, abdomen, omenta, mesenteries, and ligaments. Throughout the peritoneal cavity, numerous peritoneal folds connect organs to each other or to the abdominal wall. These folds, omenta, mesenteries, and ligaments develop from the original dorsal and ventral mesenteries, which suspend the developing gastrointestinal tract in the embryonic coolomic cavity. Some contain vessels and nerves supplying the viscera, while others help maintain the proper positioning of the viscera. Omenta. The omenta consist of two layers of peritoneum, which pass from the stomach and the first part of the duodenum to other viscera. There are two, and the greater omentum, derived from the dorsal mesentery, and the lesser omentum, derived from the ventral mesentery. Greater omentum. The greater omentum is a large apron-like peritoneal fold that attaches to the greater curvature of the stomach and the first part of the duodenum, figure 4.59. It drapes inferiorly over the transverse colon and the coils of the jejunum and ileum, see figure 4.54. Turning posteriorly, it ascends to associate with and become adherent to the peritoneum on the superior surface of the transverse colon and the anterior layer of the transverse mesocolon before arriving at the posterior abdominal wall. Usually a thin membrane, the greater omentum always contains an accumulation of fat, which may become substantial in some individuals. Additionally, there are two arteries and accompanying veins, the right and left gastro-omental vessels between this double-layered peritoneal apron just inferior to the greater curvature of the stomach, lesser omentum. The other two-layered peritoneal omentum is the lesser omentum, figure 4.60. It extends from the lesser curvature of the stomach and the first part of the duodenum to the inferior surface of the liver, figs 4.54 and 4.60. A thin membrane continuous with the peritoneal coverings of the anterior and posterior surfaces of the stomach and the first part of the duodenum. The lesser omentum is divided into a medial hepatogastric ligament, which passes between the stomach and liver, and a lateral hepatoduodenal ligament, which passes between the duodenum and liver. The hepatoduodenal ligament ends laterally as a free margin and serves as the anterior border of the omental foramen, figure 4.55. Enclosed in this free edge are the hepatic artery proper, the bile duct, and the portal vein. Additionally, the right and left gastric vessels are between the layers of the lesser omentum near the lesser curvature of the stomach. In the clinic, the greater omentum. When a laparotomy is performed and the peritoneal cavity is opened, the first structure usually encountered is the greater omentum. This fatty double-layered vascular membrane hangs like an apron from the greater curvature of the stomach, drapes over the transverse colon, and lies freely suspended within the abdominal cavity. It is often referred to as the policeman of the abdomen because of its apparent ability to migrate to any inflamed area and wrap itself around the organ to wall off inflammation. When a part of bowel becomes inflamed, it ceases peristalsis. This aperistaltic area is referred to as a local paralytic ileus. The remaining non-inflamed part of the bowel continues to move and massages the greater omentum to the region where there is no peristalsis. The localized inflammatory reaction spreads to the greater omentum, which then adheres to the diseased area of bowel. The greater omentum is also an important site for metastatic tumor spread. Direct omental spread by a transcolonic route is common for carcinoma of the ovary. As the metastases develop within the greater omentum, it becomes significantly thickened. In computed tomography imaging and during laparotomy, the thickened omentum is referred to as an omental cake. Mesenteries. Mesenteries are peritoneal folds that attach viscera to the posterior abdominal wall. They allow some movement and provide a conduit for vessels, nerves, and lymphatics to reach the viscera and include the mesentery, associated with parts of the small intestine, and the transverse mesocolon, associated with the transverse colon, and the sigmoid mesocolon, associated with the sigmoid colon. All of these are derivatives of the dorsal mesentery. The mesentery is a large fan-shaped double-layered fold of peritoneum that connects the jejunum and ileum to the posterior abdominal wall, figure 4.61. Its superior attachment is at the duodenjejunal junction just to the left of the upper lumbar part of the vertebral column and passes obliquely downward and to the right, ending at the ileocecal junction near the upper border of the right sacroiliac joint. In the fat between the two peritoneal layers of the mesentery are the arteries, veins, nerves, and lymphatics that supply the jejunum and ileum. Transverse mesocolon. The transverse mesocolon is a fold of peritoneum that connects the transverse colon to the posterior abdominal wall, figure 4.61. Its two layers of peritoneum leave the posterior abdominal wall across the interior surface of the head and body of the pancreas and pass outward to surround the transverse colon. Between its layers are the arteries, veins, nerves, and lymphatics related to the transverse colon. The anterior layer of the transverse mesocolon is adherent to the posterior layer of the greater omentum, sigmoid mesocolon. The sigmoid mesocolon is an inverted V-shaped peritoneal fold that attaches the sigmoid colon to the abdominal wall, figure 4.61. The apex of the V is near the division of the left common iliac artery into its internal and external branches, with the left limb of the descending V along the medial border of the left psoas major muscle and the right limb descending into the pelvis to end at the level of figure 4.6. On peritoneal reflections forming mesenteries outlined on the posterior abdominal wall. Vertebra C, the sigmoid and superior rectal vessels, along with the nerves and lymphatics associated with the sigmoid colon, pass through this peritoneal fold. Ligaments. Peritoneal ligaments consist of two layers of peritoneum that connect two organs to each other or attach an organ to the body wall and may form part of an omentum. They are usually named after the structures being connected. For example, the splenoidal ligament connects the left kidney to the spleen, and the gastrophrenic ligament connects the stomach to the diaphragm. Organs. Abdominal esophagus. The abdominal esophagus represents the short distal part of the esophagus located in the abdominal cavity, emerging through the right crus of the diaphragm, usually at the level of vertebra TX. It passes from the esophageal hiatus to the cardial orifice of the stomach just left of the midline, figure 4.62. Associated with the esophagus as it enters the abdominal cavity are the anterior and posterior vagal trunks, and the anterior vagal trunk consists of several smaller trunks whose fibers mostly come from the left vagus nerve. Rotation of the gut during development moves these trunks to the anterior surface of the esophagus. Similarly, the posterior vagal trunk consists of a single trunk whose fibers mostly come from the right vagus nerve, and rotational changes during development move this trunk to the posterior surface of the esophagus. Figure 4.6. 2. Abdominal esophagus. The arterial supply to the abdominal esophagus, figure 4.63, includes esophageal branches from the left gastric artery from the celiac trunk and esophageal branches from the left inferior phrenic artery from the abdominal aorta. Stomach. The stomach is the most dilated part of the gastrointestinal tract and has a J-like shape, figs 4.64 and 4.65. Positioned between the abdominal esophagus and the small intestine, the stomach is in the epigastric, umbilical, and left hypochondrium regions of the abdomen. The stomach is divided into four regions: the cardia, which surrounds the opening of the esophagus into the stomach; the fundus of the stomach, which is the area above the level of the cardial orifice; the body of the stomach, which is the largest region of the stomach; and pinch end, the pyloric part, which is divided into the pyloric antrum and pyloric canal and is the distal end of the stomach. Figure 4.63, arterial supply to the abdominal esophagus and stomach. Abdomen. The most distal portion of the pyloric part of the stomach is the pylorus, figure 4.64. It is marked on the surface of the organ by the pyloric constriction and contains a thickened ring of gastric circular muscle, the pyloric sphincter, that surrounds the distal opening of the stomach, the pyloric orifice, figs 4.64 and 4.65 billions. The pyloric orifice is just to the right of midline in a plane that passes through the lower border of vertebrae, the transpyloric plane. Other features of the stomach include the greater curvature, which is a point of attachment for the gastrosplenic ligament, and the greater omentum. The lesser curvature, which is a point of attachment for the lesser omentum, and the cardial notch, which is the superior angle created when the esophagus enters the stomach, and pontiangulus, the angular incisure, which is a bend on the lesser curvature. The arterial supply to the stomach, figure 4.63, includes the left gastric artery from the celiac trunk, the right gastric artery, often from the hepatic artery proper, pyloric antrum of stomach. Figure 4.65, radiograph using barium showing the stomach and duodenum. A, double contrast radiograph of the stomach. B, double contrast radiograph showing the duodenal cap. The right gastroomental artery from the gastroduodenal artery. The left gastroomental artery from the splenic artery end. The posterior gastric artery from the splenic artery, variant and not always present. Small intestine. The small intestine is the longest part of the gastrointestinal tract and extends from the pyloric orifice of the stomach to the ileocecal fold. This hollow tube, which is approximately 6 to 7 minutes long with a narrowing diameter from beginning to end, consists of the duodenum, the jejunum, and the ileum. Duodenum. The first part of the small intestine is the duodenum. This C-shaped structure adjacent to the head of the pancreas is 20 to 25 centimeters long and is above the level of the umbilicus. Its lumen is the widest of the small intestine, figure 4.66. It is retroperitoneal except for its beginning, which is connected to the liver by the hepatoduodenal ligament, a part of the lesser omentum. The duodenum is divided into 4 parts, figure 4.66. The superior part, first part, extends from the pyloric orifice of the stomach to the neck of the gallbladder, is just to the right of the body of vertebrae, and passes anteriorly to the bile duct, gastroduodenal artery, portal vein, and inferior vena cava. Clinically, the beginning of this part of the duodenum is referred to as the ampulla or duodenal cap, and most duodenal ulcers occur in this part of the duodenum. The descending part, second part of the duodenum, is just to the right of midline and extends from the neck of the gallbladder to the lower border of vertebrae. Its anterior surface is crossed by the transverse colon. Posterior to it is the right kidney, and medial to it is the head of the pancreas. This part of the duodenum contains the major duodenal papilla, which is the common entrance for the bile and pancreatic ducts, and the minor duodenal papilla, which is the entrance for the accessory pancreatic duct. The junction of the foregut and the midgut occurs just below the major duodenal papilla. The inferior part, third part of the duodenum, is the longest section, crossing the inferior vena cava, the aorta, and the vertebral column. In 4.66, it is crossed anteriorly by the superior mesenteric artery and vein. The ascending part, fourth part of the duodenum, passes upward on, or to the left of, the aorta to approximately the upper border of vertebrae and terminates at the duodenojejunal flexure. This duodenojejunal flexure is surrounded by a fold of peritoneum containing muscle fibers called the suspensory muscle ligament of duodenum, ligament of Treitz. The arterial supply to the duodenum, figure 4.67, includes in branches from the gastroduodenal artery and gastroduodenary from the gastroduodenary artery in duodenal branches from the anterior superior pancreaticoduodenal artery, from the gastroduodenal artery, in duodenal branches from the posterior superior pancreaticoduodenal artery, from the gastroduodenal artery, duodenal branches from the anterior inferior pancreaticoduodenal artery, from the inferior pancreaticoduodenal artery, a branch of the superior mesenteric artery, duodenal branches from the posterior inferior pancreaticoduodenal artery, from the inferior pancreaticoduodenal artery, a branch of the superior mesenteric artery, and the first jejunal branch from the superior mesenteric artery, jejunum. The jejunum and ileum make up the last two sections of the small intestine, figure 4.68. The jejunum represents the proximal 2/5. It is mostly in the left upper quadrant. Ileum of the abdomen and is larger in diameter and has a thicker wall than the ileum. Additionally, the inner mucosal lining of the jejunum is characterized by numerous prominent folds that circle the lumen plicae circularis. The less prominent arterial arcades and longer vasa recta, straight arteries, compared to those of the ileum, are a unique characteristic of the jejunum, figure 4.69. The arterial supply to the jejunum includes jejunal arteries from the superior mesenteric artery, ileum. The ileum makes up the distal 3/5 of the small intestine and is mostly in the right lower quadrant. Compared to the jejunum, the ileum has thinner walls, fewer and less prominent mucosal folds, plicae circularis, shorter vasa recta, more mesenteric fat, and more arterial arcades, figure 4.69. The ileum opens into the large intestine where the cecum and ascending colon join together. Two flaps projecting into the lumen of the large intestine, the ileocecal fold, surround the opening, figure 4.70. The flaps of the figure 4.69 differences in the arterial supply to the small intestine. A. Jejunum. B. Ileum. Figure 4.70 ileocecal junction. A. Radiograph showing ileocecal junction. B. Illustration showing ileocecal junction and the ileocecal fold. C. Endoscopic image of the ileocecal fold. Abdomen. Ileocecal fold come together at their end, forming ridges. Musculature from the ileum continues into each flap, forming a sphincter. Possible functions of the ileocecal fold include preventing reflux from the cecum to the ileum and regulating the passage of contents from the ileum to the cecum. The arterial supply to the ileum, figure 4.71, includes ileal arteries from the superior mesenteric artery and an ileal branch from the ileocolic artery from the superior mesenteric artery. In the clinic, epithelial transition between the abdominal esophagus and stomach. The gastroesophageal junction is demarcated by a transition from one epithelial type, non-keratinized stratified squamous epithelium, to another epithelial type, columnar epithelium. In some people, the histological junction does not lie at the anatomical gastroesophageal junction, but occurs more proximally in the lower third of the esophagus. This may predispose these people to esophageal ulceration and is also associated with an increased risk of adenocarcinoma. In certain conditions like gastroesophageal reflux, the stratified squamous epithelium in the esophagus can undergo metaplasia, and the epithelium in the lower esophagus is replaced by columnar epithelium, a condition called Barrett's esophagus. The presence of Barrett's esophagus predisposes these people to the development of esophageal malignancy, adenocarcinoma. In the clinic, duodenal ulceration. Duodenal ulcers usually occur in the superior part of the duodenum and are much less common than they were 50 years ago. At first, there was no treatment and patients died from hemorrhage or peritonitis. As surgical techniques developed, patients with duodenal ulcers were subjected to extensive upper gastrointestinal surgery to prevent ulcer recurrence, and for some patients the treatment was dangerous. As knowledge and understanding of the mechanisms for acid secretion in the stomach increased, Drugs were developed to block acid stimulation and secretion indirectly, histamine H2 receptor antagonists, and these have significantly reduced the morbidity and mortality rates of this disease. Pharmacological therapy can now directly inhibit the cells of the stomach that produce acid with, for example, proton pump inhibitors. Patients are also screened for bacteria Helicobacter pylori, which when eradicated by antibiotic treatment significantly reduces duodenal ulcer formation. Anatomically, duodenal ulcers tend to occur either anteriorly or posteriorly. Posterior duodenal ulcers erode either directly onto the gastroduodenal artery or, more commonly, onto the posterior superior pancreaticoduodenal artery, which can produce torrential hemorrhage, which may be fatal in some patients. Treatment may involve extensive upper abdominal surgery with ligation of the vessels or by endovascular means, whereby the radiologist may place a very fine catheter retrogradely from the femoral artery into the celiac artery. The common hepatic artery and the gastroduodenal artery are cannulated, and the bleeding area may be blocked using small coils which stem the flow of blood. Anterior duodenal ulcers erode into the peritoneal cavity, causing peritonitis. This intense inflammatory reaction and the local ileus promote adhesion of the greater omentum, which attempts to seal off the perforation. The stomach and duodenum usually contain considerable amounts of gas, which enters the peritoneal cavity and can be observed on a chest radiograph of an erect patient as subdiaphragmatic gas. In most instances, treatment for the ulcer perforation is surgical. In the clinic, examination of the upper and lower gastrointestinal tract. It is often necessary to examine the esophagus, stomach, duodenum, proximal jejunum, and colon for disease. After taking an appropriate history and examining the patient, most physicians arrange a series of simple blood tests to look for bleeding, inflammation, and tumors. The next steps in the investigation assess the three components of any loop of bowel, namely the lumen, the wall, and masses extrinsic to the bowel, which may compress or erode into it. Examination of the bowel lumen. Barium sulfate solutions may be swallowed by the patient and can be visualized using an X-ray fluoroscopy unit. The lumen can be examined for masses, e.g., polyps and tumors, and peristaltic waves can be assessed. Patients may also be given carbon dioxide releasing granules to fill the stomach so that the barium thinly coats the mucosa, resulting in images displaying fine mucosal detail. These tests are relatively simple and can be used to image the esophagus, stomach, duodenum, and small bowel. For imaging the large bowel, a barium enema can be used to introduce barium sulfate into the colon. Colonoscopy and CT colonography are also used. Examination of the bowel wall and extrinsic masses. Endoscopy is a minimally invasive diagnostic medical procedure that can be used to assess the interior surfaces of an organ by inserting a tube into the body. The instrument is typically made of a flexible plastic material through which a light source and eyepiece are attached at one end. The images are then projected to a monitor. Some systems allow passage of small instruments through the main bore of the endoscope to obtain biopsies and to also undertake small procedures, e.g. the removal of polyps. In gastrointestinal and abdominal medicine, an endoscope is used to assess the esophagus, stomach, duodenum, and proximal small bowel. 4.72 to 4.75. The tube is swallowed by the patient under light sedation and is extremely well tolerated. Assessment of the colon colonoscopy is performed by passage of the long flexible tube through the anus and into the rectum. The endoscope is then advanced into the colon to the cecum and sometimes to the terminal ileum. The patient undergoes bowel preparation before the examination to allow good visualization of the entire large bowel. Specially designed solutions are taken orally to help clear the bowel of fecal material. Air, water, and suction may be used during the examination to improve visualization. Biopsies, polyp removal, cauterization of bleeding, and stent placement can also be performed using additional instruments that can be passed through special openings in the colonoscope. Cross-sectional imaging using computed tomography or magnetic resonance is another way to assess the bowel lumen and wall. Magnetic resonance is particularly useful in assessment of the small bowel because it allows dynamic assessment of bowel distension and motility and provides good visualization of segmental or continuous bowel wall thickening in mural or mucosal ulcerations, and also can demonstrate increased vascularity of the small bowel mesentery, figure 4.7. It is usually performed in patients with inflammatory bowel diseases, such as Crohn's disease. CT colonography, also called virtual colonoscopy or CT pneumocolon, is an alternative way to visualize and assess the colon for abnormal lesions such as polyps or strictures with the use of spiral CT to produce high-resolution 3D views of the large bowel. It is less invasive than traditional colonoscopy, but to achieve good quality images, the patient needs to take bowel preparations to ensure bowel cleansing, and the colon needs to be insufflated with CO2. If a tumor is present, figure 4.77, both CT and MRI are used to assess regional disease MRI, abnormal lymph nodes MRI CT, and distant metastases CT, figure 472. The endoscope is a flexible plastic tube that can be controlled from the proximal end. Through a side portal, various devices can be inserted, which run through the endoscope and can be used to obtain biopsies and to perform minor endoluminal surgical procedures, e.g. excision of polyps. Continues, figure 4.7, 3 endoscopic images of the gastroesophageal junction. A normal, B esophageal cancer at esophageal junction, figure 4.7. 4 endoscopic image of the pyloric antrum of the stomach looking toward the pylorus. Figure 4.75 endoscopic image showing normal appearance of the second part of the duodenum. Figure 4.77 axial CT shows sigmoid colon wall thickening caused by tumor in the clinic. Meckel's diverticulum. A Meckel's diverticulum, figure 4.78, is the remnant of the proximal part of the yolk stalk vitelline duct that extends into the umbilical cord in the embryo and lies on the antimesenteric border of the ileum. It appears as a blind-ended tubular outgrowth of bowel. Although it is an uncommon finding, occurring in approximately 2% of the population, it is always important to consider the diagnosis of Meckel's diverticulum because it does produce symptoms in a small number of patients. It may contain gastric mucosa and therefore lead to ulceration and hemorrhage. Other typical complications include intussusception, diverticulitis, and obstruction. Figure 4.78, vasculature associated with a Meckel's diverticulum. A. Surgical image of Meckel's diverticulum. B. Digital subtraction angiography in the clinic. Computed tomography CT scanning and magnetic resonance imaging MRI. These imaging techniques can provide important information about the wall of the bowel that may not be obtained from barium or endoscopic studies. Thickening of the wall may indicate inflammatory change or tumor and is always regarded with suspicion. If a tumor is demonstrated, the locoregional spread can be assessed, along with lymphadenopathy and metastatic spread. Advanced imaging methods. Endoscopic ultrasound EUS uses a small ultrasound device placed on the end of the endoscope to assess the upper gastrointestinal tract. It can produce extremely high-powered views of the mucosa and submucosa and therefore show whether a tumor is resectable. It also provides guidance to the clinician when taking a biopsy in the clinic. Carcinoma of the stomach. Carcinoma of the stomach is a common gastrointestinal malignancy. Chronic gastric inflammation, gastritis, pernicious anemia, and polyps predispose the development of this aggressive cancer, which is usually not diagnosed until late in the course of the disease. Symptoms include vague epigastric pain, early fullness with eating, bleeding leading to chronic anemia and obstruction. The diagnosis may be made using barium and conventional radiology or endoscopy, which allows a biopsy to be obtained at the same time. Ultrasound scanning is used to check the liver for metastatic spread, and, if negative, computed tomography is carried out to assess for surgical resectability. If carcinoma of the stomach is diagnosed early, a curative surgical resection is possible. However, because most patients do not seek treatment until late in the disease, the overall 5-year survival rate is between 5% and 20%, with a mean survival time of between 5 and 8 months. Large intestine. The large intestine extends from the distal end of the ileum to the anus, a distance of approximately 1.5 minutes in adults. It absorbs fluids and salts from the gut contents, thus forming feces, and consists of the cecum appendix, colon, rectum, and anal canal figs. 4.7, 9, and 4.80. Beginning in the right groin as the cecum, with its associated appendix, the large intestine continues upward. As the ascending colon through the right flank and into the right hypochondrium, figure 4.81, just below the liver, it bends to the left, forming the right colic flexure, hepatic flexure, and crosses the abdomen as the transverse colon to the left hypochondrium. At this position, just below the spleen, the large intestine bends downward, forming the left colic flexure, splenic flexure, and continues as the descending colon through the left flank and into the left groin. Figure 4.80 radiograph, using barium showing the large intestine. It enters the upper part of the pelvic cavity as the sigmoid colon, continues on the posterior wall of the pelvic cavity as the rectum, and terminates as the anal canal. The general characteristics of most of the large intestine, figure 4.79, are its large internal diameter compared to that of the small intestine. Peritoneal-covered accumulations of fat, the omental appendices, are associated with the colon. The segregation of longitudinal muscle in its walls into 3 narrow bands, the taenia coli, which are primarily observed in the cecum and colon and less visible in the rectum, and the saculations of the colon, the haustra of the colon, cecum, and appendix. The cecum is the first part of the large intestine, figure 4.82. It is inferior to the ileocecal opening and in the right iliac fossa. It is generally considered to be an intraperitoneal structure because of its mobility, even though it normally is not suspended in the peritoneal cavity by a mesentery. Figure 4.8. One position of the large intestine in the 9-region organizational pattern. Figure 4.82, cecum and appendix. Abdomen. The cecum is continuous with the ascending colon at the entrance of the ileum and is usually in contact with the anterior abdominal wall. It may cross the pelvic brim to lie in the true pelvis. The appendix is attached to the posteromedial wall of the cecum, just inferior to the end of the ileum, figure 4.82. The appendix is a narrow, hollow, blind-ended tube connected to the cecum. It has large aggregations of lymphoid tissue in its walls and is suspended from the terminal ileum by the mesoappendix, figure 4.83, which contains the appendicular vessels. Its point of attachment to the cecum is consistent with the highly visible free taeniae leading directly to the base of the appendix, but the location of the rest of the appendix varies considerably, figure 4.84. It may be when posterior to the cecum or the lower ascending colon or both in a retrocecal or retrocolic position, suspended over the pelvic brim in a pelvic or descending position, and below the cecum in a subcecal location, or anterior to the terminal ileum, possibly contacting the body wall in a pre-ileal position, or posterior to the terminal ileum in a post-ileal position. The surface projection of the base of the appendix is at the junction of the lateral and middle 1/3 of a line from the anterior superior iliac spine to the umbilicus McBurney's point. People with appendicular problems may describe pain near this location. The arterial supply to the cecum and appendix, figure 4.85, includes the anterior cecal artery from the ileocolic artery, from the superior mesenteric artery, the posterior cecal artery from the ileocolic artery, from the superior mesenteric artery, and the appendicular artery from the ileocolic artery, from the superior mesenteric artery. In the clinic, appendicitis, acute appendicitis, is an abdominal emergency. It usually occurs when the appendix is obstructed by either a fecalith or enlargement of the lymphoid nodules. within the obstructed appendix, bacteria proliferate and invade the appendix wall, which becomes damaged by pressure necrosis. In some instances, this may resolve spontaneously. In other cases, inflammatory change, FIGS 4.86 and 4.87 continues and perforation ensues, which may lead to localized or generalized peritonitis. Most patients with acute appendicitis have localized tenderness in the right groin. Initially, the pain begins as a central periumbilical colicky type of pain which tends to come and go. After 6 to 10 hours, the pain tends to localize in the right iliac fossa and becomes constant. Patients may develop a fever, nausea, and vomiting. The etiology of the pain for appendicitis is described in case 1 of Chapter 1 on P48. The treatment for appendicitis is appendectomy, figure 4.87 axial CT. Shows inflamed appendix, colon. The colon extends superiorly from the cecum and consists of the ascending, transverse, descending, and sigmoid colon, figure 4.88. Its ascending and descending segments are secondarily retroperitoneal, and its transverse and sigmoid segments are intraperitoneal. At the junction of the ascending and transverse colon is the right colic flexure, which is just inferior to the right lobe of the liver, figure 4.89. A similar but more acute bend, the left colic flexure, occurs at the junction of the transverse and descending colon. This bend is just inferior to the spleen, is higher and more posterior than the right colic flexure, and is attached to the diaphragm by the phrenicocholic ligament. Immediately lateral to the ascending and descending colon are the right and left paracolic gutters, figure 4.88. These depressions are formed between the lateral margins of the ascending and descending colon and the posterolateral abdominal wall, and are gutters through which material can pass from one region of the peritoneal cavity to another, because major vessels and lymphatics are on the medial or posteromedial sides of the ascending and descending colon. A relatively blood-free mobilization of the ascending and descending colon is possible by cutting the peritoneum along these lateral paracolic gutters. The final segment of the colon, the sigmoid colon, begins above the pelvic inlet and extends to the level of vertebra C, where it is continuous with the rectum, figure 4.88. This S-shaped structure is quite mobile except at its beginning, where it continues from the descending colon, and at its end, where it continues as the rectum. Between these points, it is suspended by the sigmoid mesocolon. The arterial supply to the ascending colon, figure 4.90, includes the colic branch from the ileocolic artery, from the superior mesenteric artery, from the anterior cecal artery, from the ileocolic artery, from the superior mesenteric artery, the posterior cecal artery, from the ileocolic artery, from the superior mesenteric artery, and the right colic artery from the superior mesenteric artery. The arterial supply to the transverse colon, figure 4.90, includes the right colic artery from the superior mesenteric artery, the middle colic artery from the superior mesenteric artery, and the left colic artery from the inferior mesenteric artery. The arterial supply to the descending colon, figure 4.90, includes the left colic artery from the inferior mesenteric artery. The arterial supply to the sigmoid colon, figure 4.90, includes sigmoidal arteries from the inferior mesenteric artery. Anastomotic connections between arteries supplying the colon can result in a marginal artery that courses along the ascending, transverse, and descending parts of the large bowel, figure 4.9, rectum and anal canal. Extending from the sigmoid colon is the rectum, figure 4.91. The rectosigmoid junction is usually described as being at the level of vertebra C or at the end of the sigmoid mesocolon, because the rectum is a retroperitoneal structure. The anal canal is the continuation of the large intestine inferior to the rectum. The arterial supply to the rectum and anal canal, figure 4.92, includes the superior rectal artery from the inferior mesenteric artery, the middle rectal artery from the internal iliac artery, and the inferior rectal artery from the internal pudendal artery from the internal iliac artery. Figure 4.9 arterial supply to the rectum and anal canal. Posterior view. In the clinic, congenital disorders of the gastrointestinal tract. The normal positions of the abdominal viscera result from a complex series of rotations that the gut tube undergoes, and from the growth of the abdominal cavity to accommodate changes in the size of the developing organs. See pp. 265 to 268. A number of developmental anomalies can occur during gut development, many of which appear in the neonate or infant, and some of which are surgical emergencies. Occasionally, such disorders are diagnosed only in adults. Malrotation and midgut volvulus. Malrotation is incomplete rotation and fixation of the midgut after it has passed from the umbilical sac and returned to the abdominal colon. Figs 4.93 and 4.94. The proximal, figure 4.93, small bowel malrotation and volvulus. Radiograph of stomach, duodenum, and upper jejunum using barium. Attachment of the small bowel mesentery begins at the suspensory muscle of duodenum, ligament of Treitz, which determines the position of the duodenojejunal junction. The mesentery of the small bowel ends at the level of the ileocecal junction in the right lower quadrant. This long line of fixation of the mesentery prevents accidental twists of the gut. If the duodenojejunal flexure, or the cecum, does not end up in its usual site, the origin of the small bowel mesentery shortens, which permits twisting of the small bowel around the axis of the superior mesenteric artery. Twisting of the bowel in general is termed volvulus. Volvulus of the small bowel may lead to a reduction of blood flow and infarction. In some patients, the cecum ends up in the midabdomen. From the cecum and the right side of the colon, a series of peritoneal folds, Ladd's bands, develop that extend to the right undersurface of the liver and compress the duodenum. A small bowel volvulus may then occur, as well as duodenal obstruction. Emergency surgery may be necessary to divide the bands. Figure 4.94, small bowel malrotation. Radiograph of stomach, duodenum, and jejunum using barium. In the clinic, bowel obstruction. A bowel obstruction can be either functional or due to a true obstruction. Mechanical obstruction is caused by an intraluminal, mural, or extrinsic mass, which can be secondary to a foreign body, obstructing tumor in the wall, or extrinsic compression from an adhesion or embryological band. Figure 4.95. A functional obstruction is usually due to an inability of the bowel to peristalse, which again has a number of causes, and most frequently is a post-surgical state due to excessive intraoperative bowel handling. Other causes may well include abnormality of electrolytes, e.g. sodium and potassium, rendering the bowel paralyzed until correction has occurred. The signs and symptoms of obstruction depend on the level at which the obstruction has occurred. The primary symptom is central abdominal, intermittent colicky pain, as the peristaltic waves try to overcome the obstruction. Abdominal distension will occur if it is a low obstruction distal, allowing more proximal loops of bowel to fill with. Plicae circularis, figure 4.95. This radiograph of the abdomen, antero-posterior view, demonstrates a number of dilated loops of small bowel. Small bowel can be identified by the plicae circularis that pass from wall to wall as indicated. The large bowel is not dilated. The cause of the small bowel dilatation is an adhesion after pelvic surgery. Fluid. A high obstruction in the proximal small bowel may not produce abdominal distension. Vomiting and absolute constipation, including the inability to pass flatus, will ensue. Early diagnosis is important because considerable fluid and electrolytes enter the bowel lumen and fail to be reabsorbed, which produces dehydration and electrolyte abnormalities. Furthermore, the bowel continues to distend, compromising the blood supply within the bowel wall, which may lead to ischemia and perforation. The symptoms and signs are variable and depend on the level of obstruction. Small bowel obstruction is typically caused by adhesions following previous surgery, and history should always be sought for any operations or abdominal interventions, e.g., previous appendectomy. Other causes include bowel passing into hernias, e.g., inguinal, and bowel twisting on its own mesentery volvulus. Examination of hernia orifices is mandatory in patients with bowel obstruction. Figure 4.96, Figure 4.96 coronal CT demonstrates dilated and fluid-filled loops of small bowel in patient with small bowel obstruction. In the clinic, large bowel obstruction is commonly caused by a tumor. Other potential causes include hernias and inflammatory diverticular disease of the sigmoid colon. Figure 4.97. The treatment is intravenous replacement of fluid and electrolytes, analgesia, and relief of obstruction. The passage of a nasogastric tube allows aspiration of fluid from the Figure 4.97 coronal CT of abdomen shows fluid-filled and dilated ascending and transverse colon in patient with large bowel obstruction. Stomach. In many instances, small bowel obstruction, typically secondary to adhesions, will settle with non-operative management. Large bowel obstruction may require an urgent operation to remove the obstructing lesion, or a temporary bypass procedure, e.g., defunctioning colostomy. Figure 4.98. Figure 4.98. This oblique radiograph demonstrates contrast passing through a colonic stent that has been placed to relieve bowel obstruction prior to surgery. In the clinic, diverticular disease. Diverticular disease is the development of multiple colonic diverticula, predominantly throughout the sigmoid colon, though the whole colon may be affected. Figure 4.99. The sigmoid colon has the smallest diameter of any portion of the colon and is therefore the site where intraluminal pressure is potentially the highest. Poor dietary fiber intake and obesity are also linked to diverticular disease. The presence of multiple diverticula does not necessarily mean the patient requires any treatment. Moreover, many patients have no other symptoms or signs. Descending colon, Figure 4.99. This double contrast barium enema demonstrates numerous small outpouchings throughout the distal large bowel, predominantly within the descending colon and the sigmoid colon. These Moreover, many patients have no other symptoms or signs. Descending colon, Figure 4.99. This double contrast barium enema demonstrates numerous small outpouchings throughout the distal large bowel, predominantly within the descending colon and the sigmoid colon. These small outpouchings are diverticula and in most instances remain quiescent. Patients tend to develop symptoms and signs when the neck of the diverticulum becomes obstructed by feces and becomes infected. Inflammation may spread along the wall, causing abdominal pain. When the sigmoid colon becomes inflamed, diverticulitis, abdominal pain, and fever ensue. Figure 4.100. Because of the anatomical position of the sigmoid colon, there are a number of complications that may occur. The diverticula can perforate to form an abscess in the pelvis. The inflammation may produce an inflammatory mass obstructing the left ureter. Inflammation may also spread to the bladder, producing a fistula between the sigmoid colon and the bladder. In these circumstances, patients may develop a urinary tract infection and rarely have fecal material and gas passing per urethra. The diagnosis is based upon clinical examination and often CT scanning. In the first instance, patients will be treated with antibiotic therapy, however. A surgical resection may be necessary if symptoms persist. Figure 4.100 axial CT of inflamed sigmoid colon in patient with diverticulitis. In the clinic, ostomies. It is occasionally necessary to surgically externalize bowel to the anterior abdominal wall. Externalization of bowel plays an important role in patient management. These extra-anatomical bypass procedures use our anatomical knowledge and in many instances are life-saving. Gastrostomy is performed when the stomach is attached to the anterior abdominal wall, and a tube is placed through the skin into the stomach. Typically, this is performed to feed the patient when it is impossible to take food and fluid orally, e.g. complex head and neck cancer. The procedure can be performed either surgically or through a direct needle stick puncture under sedation in the anterior abdominal wall. Jejunostomy. Similarly, the jejunum is brought to the anterior abdominal wall and fixed. The jejunostomy is used as a site where a feeding tube is placed through the anterior abdominal wall into the proximal efferent small bowel. Ileostomy. An ileostomy is performed when small bowel contents need to be diverted from the distal bowel. An ileostomy is often performed to protect a distal surgical anastomosis, such as in the colon, to allow healing after surgery. Colostomy. There are a number of instances when a colostomy may be necessary. In many circumstances, it is performed to protect the distal large bowel after surgery. A further indication would include large bowel obstruction with imminent perforation, wherein a colostomy allows decompression of the bowel and its contents. This is a safe and temporizing procedure performed when the patient is too unwell for extensive bowel surgery. It is relatively straightforward and carries reduced risk, preventing significant morbidity and mortality. An end colostomy is necessary when the patient has undergone a surgical resection of the rectum and anus, typically for cancer. Ileal conduit. An ileal conduit is an extra-anatomical procedure and is performed after resection of the bladder for tumor. In this situation, a short segment of small bowel is identified. The bowel is divided twice to produce a 20 cm segment of small bowel on its own mesentery. This isolated segment of bowel is used as a conduit. The remaining bowel is joined together. The proximal end is anastomosed to the ureters, and the distal end is anastomosed to the anterior abdominal wall. Hence, urine passes from the kidneys into the ureters and through the short segment of small bowel to the anterior abdominal wall. When patients have either an ileostomy, colostomy, or ileal conduit, it is necessary for them to fix a collecting bag onto the anterior abdominal wall. Contrary to one's initial thoughts, these bags are tolerated extremely well by most patients and allow patients to live a nearly normal and healthy life. Liver. The liver is the largest visceral organ in the body and is primarily in the right hypochondrium and epigastric region, extending into the left hypochondrium, or in the right upper quadrant, extending into the left upper quadrant. Figure 4.11. Surfaces of the liver include a diaphragmatic surface in the anterior, superior, and posterior directions, and a visceral surface in the inferior direction. Figure 4.1. A visual diaphragmatic surface. The diaphragmatic surface of the liver, which is smooth and domed, lies against the inferior surface of the diaphragm. Figure 4.103. Associated with it are the subphrenic and hepatorenal recesses. Figure 4.12. The subphrenic recess separates the diaphragmatic surface of the liver from the diaphragm and is divided into right and left areas by the falciform ligament, a structure derived from the ventral mesentery in the embryo. The hepatorenal recess is a part of the peritoneal cavity on the right side between the liver and the right kidney and right suprarenal gland. The subphrenic and hepatorenal recesses are continuous anteriorly. Liver, visceral surface. The visceral surface of the liver is covered with visceral peritoneum except in the fossa for the gallbladder and at the porta hepatis gateway to the liver. Figure 4.104. And structures related to it include the following. Figure 4.105. Esophagus. Inserts in right anterior part of the stomach and superior part of the duodenum. Lesser omentum. It's in gallbladder. Right colic flexure, insert right transverse colon, right kidney, and in right suprarenal gland. The porta hepatis serves as the point of entry into the liver for the hepatic arteries and the portal vein, and the exit point for the hepatic ducts. Figure 4.104. Associated ligaments. The liver is attached to the anterior abdominal wall by the falciform ligament and, except for a small area of the figure 4.104 visceral surface of the liver, A. Illustration: B. Abdominal computed tomogram with contrast in the axial plane. Abdomen, liver against the diaphragm, the bare area. The liver is almost completely surrounded by visceral peritoneum, figure 4.105. Additional folds of peritoneum connect the liver to the stomach, hepatogastric ligament, the duodenum hepatoduodenal ligament, and the diaphragm, right and left triangular ligaments, and anterior and posterior coronary ligaments. The bare area of the liver is a part of the liver on the diaphragmatic surface, where there is no intervening peritoneum between the liver and the diaphragm, figure 4.105. The interior boundary of the bare area is indicated by a reflection of peritoneum, the anterior coronary ligament, while in the posterior boundary of the bare area is indicated by a reflection of peritoneum, the posterior coronary ligament. Where the coronary ligaments come together laterally, they form the right and left triangular ligaments. Lobes. The liver is divided into right and left lobes by the falciform ligament anterosuperiorly, and the fissure for the ligamentum venosum and ligamentum teres on the visceral surface, figure 4.104. The right lobe of the liver is the largest lobe, whereas the left lobe of the liver is smaller. The quadrate and caudate lobes are described as arising from the right lobe of the liver, but functionally are distinct. And quadrate lobe is visible on the anterior part of the visceral surface of the liver and is bounded on the left by the fissure for the ligamentum teres and on the right by the fossa for the gallbladder. Functionally, it is related to the left lobe of the liver. The caudate lobe is visible on the posterior part of the visceral surface of the liver. It is bounded on the left by the fissure for the ligamentum venosum and on the right by the groove for the inferior vena cava. Functionally, it is separate from the right and the left lobes of the liver. The arterial supply to the liver includes the right hepatic artery from the hepatic artery proper, a branch of the common hepatic artery from the celiac trunk, and the left hepatic artery from the hepatic artery proper, a branch of the common hepatic artery from the celiac trunk. Gallbladder. The gallbladder is a pear-shaped sac lying on the visceral surface of the right lobe of the liver in a fossa between the right and quadrate lobes, figure 4.1. It has a rounded end fundus of the gallbladder, which may project from the inferior border of the liver in a 330 figure 4.105 posterior view of the bare area of the liver and associated ligaments. A major part in the fossa, body of the gallbladder, which may be against the transverse colon and the superior part of the duodenum, and a narrow part, neck of the gallbladder with mucosal folds forming the spiral fold. The arterial supply to the gallbladder, figure 4.106, is the cystic artery from the right hepatic artery, a branch of the hepatic artery proper. The gallbladder receives, concentrates, and stores bile from the liver. Pancreas. The pancreas lies mostly posterior to the stomach figs, 4.107 and 4.108. It extends across the posterior abdominal wall from the duodenum on the right to the spleen on the left. The pancreas is secondarily retroperitoneal except for a small part of its tail and consists of a head, uncinate process, neck, body, and tail. And the head of the pancreas lies within the C-shaped concavity of the duodenum. Abdomen. Projecting from the lower part of the head is the uncinate process, which passes posterior to the superior mesenteric vessels, and the neck of the pancreas is anterior to the superior mesenteric vessels, posterior to the neck of the pancreas. The superior mesenteric and splenic veins join to form the portal vein. The body of the pancreas is elongate and extends from the neck to the tail of the pancreas. The tail of the pancreas passes between layers of the splenorenal ligament. The pancreatic duct begins in the tail of the pancreas, figure 4.109. It passes to the right through the body of the pancreas, and after entering the head of the pancreas turns inferiorly. In the lower part of the head of the pancreas, the pancreatic duct joins the bile duct. The joining of these two structures forms the hepatopancreatic ampulla of Vater, which enters the descending second part of the duodenum at the major duodenal papilla. Surrounding the ampulla is the sphincter of Oddi, which is a collection of smooth muscles. The accessory pancreatic duct empties into the duodenum just above the major duodenal papilla at the minor duodenal papilla, figure 4.109. If the accessory duct is followed from the minor papilla into the head of the pancreas, a branch point is discovered. One branch continues to the left through the head of the pancreas and may connect with the pancreatic duct at the point where it turns inferiorly. And a second branch descends into the lower part of the head of the pancreas, anterior to the pancreatic duct, and ends in the uncinate process. The main and accessory pancreatic ducts usually communicate with each other. The presence of these two ducts reflects the embryological origin of the pancreas from dorsal and ventral buds from the foregut. The arterial supply to the pancreas, figure 4.110, includes the gastroduodenal artery from the common hepatic artery, a branch of the celiac trunk, anterior superior pancreaticoduodenal artery from the gastroduodenal artery, and posterior superior pancreaticoduodenal artery from the gastroduodenal artery, sand and dorsal pancreatic artery from the inferior pancreatic artery, a branch of the splenic artery, great pancreatic artery from the inferior pancreatic artery, a branch of the splenic artery, inferior pancreaticoduodenal artery from the inferior pancreaticoduodenal artery, a branch of the superior mesenteric artery, and posterior inferior pancreaticoduodenal artery from the inferior pancreaticoduodenal artery, a branch of the superior mesenteric artery. In the clinic, annular pancreas. The pancreas develops from ventral and dorsal buds from the foregut. The dorsal bud forms most of the head, neck, and body of the pancreas. The ventral bud rotates around the bile duct to form part of the head in the uncinate process. If the ventral bud splits becomes bifid, the two segments may encircle the duodenum. The duodenum is therefore constricted and may even undergo atresia and be absent at birth because of developmental problems. After birth, the child may fail to thrive and may vomit due to poor gastric emptying. Sometimes an annular pancreas is diagnosed in utero by ultrasound scanning. The obstruction of the duodenum may prevent the fetus from swallowing enough amniotic fluid, which may increase the overall volume of amniotic fluid in the amniotic sac surrounding the fetus polyhydramnios. In the clinic, pancreatic cancer. Pancreatic cancer accounts for a significant number of deaths and is often referred to as the silent killer. Malignant tumors of the pancreas may occur anywhere within the pancreas, but are most frequent within the head and the neck. There are a number of nonspecific findings in patients with pancreatic cancer, including upper abdominal pain, loss of appetite, and weight loss. Depending on the exact site of the cancer, obstruction of the bile duct may occur, which can produce obstructive jaundice. Although surgery is indicated in patients where there is a possibility of cure, most detected cancers have typically spread locally, invading the portal vein and superior mesenteric vessels, and may extend into the porta hepatis. Lymph node spread also is common, and these factors would preclude curative surgery. Given the position of the pancreas, a surgical resection is a complex procedure involving resection of the region of pancreatic tumor, usually with part of the duodenum, necessitating a complex bypass procedure. Duct system for bile. The duct system for the passage of bile extends from the liver, connects with the gallbladder, and empties into the descending part of the duodenum, figure 4.1. The coalescence of ducts begins in the liver parenchyma and continues until the right and left hepatic ducts are formed. These drain the respective lobes of the liver. The two hepatic ducts combine to form the common hepatic duct, which runs near the liver, with the hepatic artery proper and portal vein in the free margin of the lesser omentum. As the common hepatic duct continues to descend, it is joined by the cystic duct from the gallbladder. This completes the formation of the bile duct. At this point, the bile duct lies to the right of the hepatic artery proper, and usually to the right of and anterior to the portal vein in the free margin of the lesser omentum. The omental foramen is posterior to these structures at this point. The bile duct continues to descend, passing posteriorly to the superior part of the duodenum before joining with the pancreatic duct to enter the descending part of the duodenum at the major duodenal papilla. Figure 4.111. Figure 4.11 bile drainage. A. Duct system for passage of bile. B. Percutaneous transhepatic cholangiogram demonstrating the bile duct system. Spleen. The spleen develops as part of the vascular system in the part of the dorsomesentery that suspends the developing stomach from the body wall. In the adult, the spleen lies against the diaphragm in the area of rib 9 to rib X, figure 4.112. It is therefore in the left upper quadrant or left hypochondrium of the abdomen. The spleen is connected to the greater curvature of the stomach by the gastrosplenic ligament, which contains the short gastric and gastromental vessels, and left kidney by the splenorenal ligament, figure 4.113, which contains the splenic vessels. Both these ligaments are parts of the greater omentum. The spleen is surrounded by visceral peritoneum, except in the area of the hilum on the medial surface of the spleen, figure 4.114. The splenic hilum is the entry point for the splenic vessels, and occasionally the tail of the pancreas reaches this area. The arterial supply to the spleen, figure 4.115, is the splenic artery from the celiac trunk, figure 4.112 spleen. Arterial supply to the spleen in the clinic, segmental anatomy of the liver. For many years, the segmental anatomy of the liver was of little importance. However, since the development of liver resection surgery, the size, shape, and segmental anatomy of the liver have become clinically important, especially with regard to liver resection for metastatic disease. Indeed, with detailed knowledge of the segments, curative surgery can be performed in patients with tumor metastases. The liver is divided by the principal plane, which divides the organ into halves of approximately equal size. This imaginary line is defined by a parasagittal line that passes through the gallbladder fossa to the inferior vena cava. It is in this plane that the middle hepatic vein is found. Importantly, the principal plane divides the left half of the liver from the right half. The lobes of the liver are unequal in size and bear only little relevance to operative anatomy in the clinic. Kant. The traditional 8-segment anatomy of the liver relates to the hepatic arterial portal and biliary drainage of these segments, figure 4.116. The caudate lobe is defined as segment Y, and the remaining segments are numbered in a clockwise fashion up to segment 8. The features are extremely consistent between individuals. From a surgical perspective, a right hepatectomy would involve division of the liver in the principal plane in which segments V, 7, and 7 would be removed, leaving segments I, 2, 2, and 4th in the clinic. Gallstones. Gallstones are present in approximately 10% of people over the age of 40 and are more common in women. They consist of a variety of components, but are predominantly a mixture of cholesterol and bile pigment. They may undergo calcification, which can be demonstrated on plain radiographs. Gallstones may be visualized incidentally as part of a routine abdominal ultrasound scan, figure 4.117, or on a plain radiograph. The easiest way to confirm the presence of gallstones is by performing a fasting ultrasound examination of the gallbladder. The patient refrains from eating for 6 hours to ensure the gallbladder is well distended, and there is little shadowing from overlying bowel gas. The examination may also identify bile duct dilation and the presence of cholecystitis. Magnetic resonance cholangiopancreatography, MRCP, is another way to image the gallbladder and biliary tree. MRCP uses fluid present in the bile ducts and in the pancreatic duct as a contrast agent to show stones as well as filling defects within the gallbladder and intrahepatic or extrahepatic bile ducts. It can demonstrate strictures in the biliary tree and can also be used to visualize liver and pancreatic anatomy, figure 4.118. From time to time, gallstones impact in the region of Hartmann's pouch, which is a bulbous region of the neck of the gallbladder. When the gallstone lodges in this area, the gallbladder cannot empty normally, and contractions of the gallbladder wall produce severe pain. If this persists, a figure 4.117 gallbladder containing multiple stones, ultrasound scan, cholecystectomy, removal of the gallbladder may be necessary. Sometimes the gallbladder may become inflamed cholecystitis. If the inflammation involves the related parietal peritoneum of the diaphragm, pain may not only occur in the right upper quadrant of the abdomen, but may also be referred to the shoulder on the right side. This referred pain is due to the innervation of the visceral peritoneum of the diaphragm by spinal cord levels C3 to C5 that also innervate skin over the shoulder. In this case, one somatic sensory region of low sensory output diaphragm is referred to another somatic sensory region of high sensory output dermatomes. From time to time, small gallstones pass into the bile duct and are trapped in the region of the sphincter of the ampulla, which obstructs the flow of bile into the duodenum. This in turn produces jaundice, ERCP. Endoscopic retrograde cholangiopancreatography, ERCP, can be undertaken to remove obstructing gallstones within the biliary tree. This procedure combines endoluminal endoscopy with fluoroscopy to diagnose and treat problems in the biliary endoscopic ERCP. This in turn, from time to time, small gallstones pass into the bile duct and are trapped in the region of the sphincter of the ampulla, which obstructs the flow of bile into the duodenum. This in turn produces jaundice, ERCP. Endoscopic retrograde cholangiopancreatography, ERCP, can be undertaken to remove obstructing gallstones within the biliary tree. This procedure combines endoluminal endoscopy with fluoroscopy to diagnose and treat problems in the biliary and pancreatic ducts. An endoscope with a side-viewing optical system is advanced through the figure 4.18 magnetic resonance cholangiopancreatography, MRCP, in the coronal plane. Esophagus and stomach, and placed in the second part of the duodenum, where the major papilla, the ampulla of Vater, is identified. This is where the pancreatic duct converges with the common bile duct. The papilla is initially examined for possible abnormalities, stuck stone, or malignant growth, and a biopsy may be taken if necessary. Then either the bile duct or pancreatic duct is cannulated, and a small amount of radiopaque contrast medium is injected to visualize either the bile duct cholangiogram or pancreatic duct pancreatogram, figure 4.119. If a stone is present, it can be removed with a stone basket or an extraction balloon. Usually, a sphincterotomy is performed before stone removal to ease its passage through the distal bile duct. In cases of biliary tree obstruction caused by benign or malignant strictures, a stent can be placed into the common bile duct or into one of the main hepatic ducts to allow opening of the narrowed segment. The patency of the newly inserted stent is confirmed by installation of more contrast medium to demonstrate free flow of contrast through the stent. Fig 4.19 endoscopic retrograde cholangiopancreatography ARCP of biliary system. In the clinic, jaundice. Jaundice is a yellow discoloration of the skin caused by excess bile pigment bilirubin within the plasma. The yellow color is best appreciated by looking at the normally white sclerae of the eyes, which turn yellow. The extent of the elevation of the bile pigments and the duration for which they have been elevated account for the severity of jaundice. Simplified explanation to understanding the types of jaundice and their anatomical causes. When red blood cells are destroyed by the reticuloendothelial system, the iron from the hemoglobin molecule is recycled, whereas the porphyrin ring globin compounds are broken down to form fat-soluble bilirubin. On reaching the liver via the bloodstream, the fat-soluble bilirubin is converted to a water-soluble form of bilirubin. This water-soluble bilirubin is secreted into the biliary tree. In the clinic, spleen disorders. From a clinical point of view, there are two main categories of spleen disorders: rupture and enlargement. Splenic rupture. This tends to occur when there is localized trauma to the left upper quadrant. It may be associated with left lower rib fractures. Because the spleen has such an extremely thin capsule, it is susceptible to injury even when there is no damage to surrounding structures, and because the spleen is highly vascular, when ruptured, it bleeds profusely into the peritoneal cavity. Splenic rupture should always be suspected with blunt abdominal injury. Current treatments preserve as much of the spleen as possible, but some patients require splenectomy. Splenic enlargement. The spleen is an organ of the reticuloendothelial system involved in hematopoiesis and immunological surveillance. Diseases that affect the reticuloendothelial system, e.g. leukemia or lymphoma, may produce generalized lymphadenopathy and enlargement of the spleen, splenomegaly, figure 4.120. The spleen often enlarges when performing its normal physiological functions, such as when clearing microorganisms and particulates from the circulation, producing increased antibodies in the course of sepsis, or removing deficient or destroyed erythrocytes, e.g. in thalassemia and spherocytosis. Splenomegaly may also be a result of increased venous pressure caused by congestive heart failure, splenic vein thrombosis, or portal hypertension. An enlarged spleen is prone to rupture and then in turn into the bowel, where it forms the dark color of the stool. Prehepatic jaundice. This type of jaundice is usually produced by conditions where there is an excessive breakdown of red blood cells, e.g. in incompatible blood transfusion and hemolytic anemia. Hepatic jaundice. The complex biochemical reactions for converting fat-soluble into water-soluble bilirubin may be affected by inflammatory change within the liver, e.g. from hepatitis or chronic liver disease such as liver cirrhosis, and poisons, e.g. paracetamol overdose. Posthepatic jaundice. Any obstruction of the biliary tree can produce jaundice, but the two most common causes are gallstones within the bile duct and an obstructing tumor at the head of the pancreas. Fig. 412, coronal CT of the abdomen containing a massively enlarged spleen, splenomegaly. Arterial supply. The abdominal aorta begins at the aortic hiatus of the diaphragm, anterior to the lower border of vertebra texii at figure 4.121. It descends through the abdomen, anterior to the vertebral bodies, and by the time it ends at the level of vertebra live, it is slightly to the left of midline. The terminal branches of the abdominal aorta are the two common iliac arteries. Anterior branches of the abdominal aorta. The abdominal aorta has anterior, lateral, and posterior branches as it passes through the abdominal cavity. The three anterior branches supply the gastrointestinal viscera, the celiac trunk, and the superior mesenteric and inferior mesenteric arteries, figure 4.121. The primitive gut tube can be divided into foregut, midgut, and hindgut regions. The boundaries of these, figure 4.12. Anterior branches of the abdominal aorta, abdomen. Regions are directly related to the areas of distribution of the three anterior branches of the abdominal aorta, figure 4.122. The foregut begins with the abdominal esophagus and ends just inferior to the major duodenal papilla, midway along the descending part of the duodenum. It includes the abdominal esophagus, stomach, figure 4.12, two divisions of the gastrointestinal tract into foregut, midgut, and hindgut, summarizing the primary arterial supply to each segment: duodenum, superior to the major papilla, liver, pancreas, and gallbladder. The spleen also develops in relation to the foregut region. The foregut is supplied by the celiac trunk. The midgut begins just inferior to the major duodenal papilla in the descending part of the duodenum and ends at the junction between the proximal 2/3 and distal 1/3 of the transverse colon. It includes the duodenum inferior to the major duodenal papilla, jejunum, ileum, cecum, appendix, ascending colon, and right 2/3 of the transverse colon. The midgut is supplied by the superior mesenteric artery, figure 4.122. The hindgut begins just before the left colic flexure, the junction between the proximal 2/3 and distal 1/3 of the transverse colon, and ends midway through the anal canal. It includes the left 1/3 of the transverse colon, descending colon, sigmoid colon, rectum, and upper part of the anal canal. The hindgut is supplied by the inferior mesenteric artery, figure 4.122, celiac trunk. The celiac trunk is the anterior branch of the abdominal aorta supplying the foregut. It arises from the abdominal aorta immediately below the aortic hiatus of the diaphragm, figure 4.123, anterior to the upper part of vertebrae. It immediately divides into the left gastric, splenic, and common hepatic arteries. Left gastric artery. The left gastric artery is the smallest branch of the celiac trunk. It ascends to the cardioesophageal junction and sends esophageal branches upward to the abdominal part of the esophagus, figure 4.123. Some of these branches continue through the esophageal hiatus of the diaphragm and anastomos, with esophageal branches from the thoracic aorta. The left gastric artery itself turns to the right and descends along the lesser curvature of the stomach in the lesser omentum. It supplies both surfaces of the stomach in this area and anastomoses with the right gastric artery, abdomen, splenic artery. The splenic artery, the largest branch of the celiac trunk, takes a tortuous course to the left along the superior border of the pancreas, figure 4.12. It travels in the splenorenal ligament and divides into numerous branches, which enter the hilum of the spleen. As the splenic artery passes along the superior border of the pancreas, it gives off numerous small branches to supply the neck, body, and tail of the pancreas. Figure 4. Approaching the spleen, the splenic artery gives off short gastric arteries, which pass through the gastrosplenic ligament to supply the fundus of the stomach. It also gives off the left gastroomental artery, which runs to the right along the greater curvature of the stomach, and anastomoses with the right gastroomental artery, common hepatic artery. The common hepatic artery is a medium-sized branch of the celiac trunk that runs to the right and divides into its two terminal branches, the hepatic artery proper and the gastroduodenal artery, figs 4.123 and 4.124. The hepatic artery proper ascends toward the liver in the free edge of the lesser omentum. It runs to the left of the bile duct and anterior to the portal vein, and divides into the right and left hepatic arteries near the porta hepatis, figure 4.125. As the right hepatic artery nears the liver, it gives off the cystic artery to the gallbladder. The right gastric artery often originates from the hepatic artery proper, but it can also arise from the common hepatic artery or from the left hepatic, gastroduodenal, or supraduodenal arteries. It courses to the left and descends along the lesser curvature of the stomach in the lesser omentum, supplies adjacent areas of the stomach, and anastomoses with the left gastric artery. The gastroduodenal artery may give off the supraduodenal artery and does give off the posterior superior pancreaticoduodenal artery near the upper border of the superior part of the duodenum. After these branch, the gastroduodenal artery continues descending posterior to the superior part of the duodenum, reaching the lower border of the superior part of the duodenum. The gastroduodenal artery divides into its terminal branches, the right gastromental artery and the anterior superior pancreaticoduodenal artery. Figure 4.124. The right gastroomental artery passes to the left along the greater curvature of the stomach, eventually anastomosing with the left gastroomental artery from the splenic artery. The right gastroomental artery sends branches to both surfaces of the stomach, and additional branches descend into the greater omentum. The anterior superior pancreaticoduodenal artery descends and, along with the posterior superior pancreaticoduodenal artery, supplies the head of the pancreas and the duodenum. Figure 4.124. These vessels eventually anastomose with the anterior and posterior branches of the inferior pancreaticoduodenal artery. Figure 4.12. 5. Distribution of the common hepatic artery. Superior mesenteric artery. The superior mesenteric artery is the anterior branch of the abdominal aorta supplying the midgut. It arises from the abdominal aorta immediately below the celiac artery, figure 4.126, anterior to the lower part of vertebra Lee. The superior mesenteric artery is crossed anteriorly by the splenic vein in the neck of the pancreas. Posterior to the artery are the left renal vein, the uncinate process of the pancreas, and the inferior part of the duodenum. After giving off its first branch, the inferior pancreaticoduodenal artery, the superior mesenteric artery gives off jejunal and ileal arteries on its left, figure 4.126, branching from the right side of the main trunk of the superior mesenteric artery are 3 vessels: the middle colic, right colic, and ileocolic arteries, which supply the terminal ileum, cecum, ascending colon, and 2/3 of the transverse colon. Inferior pancreaticoduodenal artery. The inferior pancreaticoduodenal artery is the first branch of the superior mesenteric artery. It divides immediately into anterior and posterior branches, which ascend on the corresponding sides of the head of the pancreas. Superiorly, these arteries anastomose with anterior and posterior superior pancreaticoduodenal arteries. See figs 4.125 and 4.126. This arterial network supplies the head and uncinate process of the pancreas and the duodenum. Jejunal and ileal arteries. Distal to the inferior pancreaticoduodenal artery, the superior mesenteric artery gives off numerous branches. Arising on the left is a large number of jejunal and ileal arteries supplying the jejunum and most of the ileum, figure 4.127. These branches leave the main trunk of the artery, pass between 2 layers of the mesentery, and form anastomosing arches or arcades as they pass outward to supply the small intestine. The number of arterial arcades increases distally along the gut. There may be single and then double arcades in the area of the jejunum with a continued increase in the number. Figure 4.127, superior mesenteric artery. A. Distribution of the superior mesenteric artery. B. Digital subtraction angiography of the superior mesenteric artery and its branches. Of arcades moving into and through the area of the ileum. Extending from the terminal arcade are vasa recta straight arteries, which provide the final direct vascular supply to the walls of the small intestine. The vasa recta supplying the jejunum are usually long and close together, forming narrow windows visible in the mesentery. The vasa recta supplying the ileum are generally short and far apart, forming low, broad windows. Middle colic artery. The middle colic artery is the first of the 3 branches from the right side of the main trunk of the superior mesenteric artery. Figure 4.127. Arising as the superior mesenteric artery emerges from beneath the pancreas, the middle colic artery enters the transverse mesocolon and divides into right and left branches. the right branch anastomosis with the right colic artery, while the left branch anastomosis with the left colic artery, which is a branch of the inferior mesenteric artery, right colic artery. Continuing distally along the main trunk of the superior mesenteric artery, the right colic artery is the second of the three branches from the right side of the main trunk of the superior mesenteric artery. Figure 4.126. It is an inconsistent branch and passes to the right in a retroperitoneal position to supply the ascending colon. Nearing the colon, it divides into a descending branch, which anastomoses with the ileocolic artery, and an ascending branch, which anastomoses with the middle colic artery, ileocolic artery. The final branch arising from the right side of the superior mesenteric artery is the ileocolic artery, figure 4.127. This passes downward and to the right toward the right iliac fossa, where it divides into superior and inferior branches. And the superior branch passes upward along the ascending colon to anastomose with the right colic artery. The inferior branch continues toward the ileocolic junction, dividing into colic, cecal, appendicular, and ileo branches, figure 4.127. The specific pattern of distribution and origin of these branches is variable. Concolic branch crosses to the ascending colon and passes upward to supply the first part of the ascending colon. Anterior and posterior cecal branches, arising either as a common trunk or as separate branches, supply corresponding sides of the cecum. The appendicular branch enters the free margin of and supplies the mesoappendix and the appendix. The ileoleo branch passes to the left and ascends to supply the final part of the ileum before anastomosing with the superior mesenteric artery, inferior mesenteric artery. The inferior mesenteric artery is the anterior branch of the abdominal aorta that supplies the hindgut. It is the smallest of the three anterior branches of the abdominal aorta and arises anterior to the body of vertebrae. Initially, the inferior mesenteric artery descends anteriorly to the aorta and then passes to the left as it continues inferiorly, figure 4.128. Its branches include the left colic artery, several sigmoid arteries, and the superior rectal artery. Left colic artery. A left colic artery is the first branch of the inferior mesenteric artery, figure 4.128. It ascends retroperitoneally, dividing into ascending and descending branches. And the ascending branch passes anteriorly to the left kidney, then enters the transverse mesocolon and passes superiorly to supply the upper part of the descending colon and the distal part of the transverse colon. It anastomoses with branches of the middle colic artery. The descending branch passes inferiorly, supplying the lower part of the descending colon, and anastomoses with the first sigmoid artery. Sigmoid arteries. The sigmoid arteries consist of 2 to 4 branches which descend to the left in the sigmoid mesocolon to supply the lowest part of the descending colon and the sigmoid colon, figure 4.128. These branches anastomose superiorly with branches from the left colic artery and inferiorly with branches from the superior rectal artery. Superior rectal artery. The terminal branch of the inferior mesenteric artery is the superior rectal artery, figure 4.128. This vessel descends into the pelvic cavity in the sigmoid mesocolon, crossing the left common iliac vessels. Opposite vertebra C, the superior rectal artery divides. The 2 terminal branches descend on each side of the rectum, dividing into smaller branches in the wall of the rectum. These smaller branches continue inferiorly to the level of the internal anal sphincter, anastomosing along the way with branches from the middle rectal arteries, from the internal iliac artery, and the inferior rectal arteries from the internal pudendal artery. Fig. 4.128 Inferior mesenteric artery. A. Distribution of the inferior mesenteric artery. B. Digital subtraction angiography of the inferior mesenteric artery and its branches in the clinic. Vascular supply to the gastrointestinal system. The abdominal parts of the gastrointestinal system are supplied mainly by the celiac trunk and the superior mesenteric and inferior mesenteric arteries. Figure 4.129. The celiac trunk supplies the lower esophagus, stomach, superior part of the duodenum, and proximal half of the descending part of the duodenum. The superior mesenteric artery supplies the rest of the duodenum, the jejunum, the ileum, the ascending colon, and the proximal 2/3 of the transverse colon. The inferior mesenteric artery supplies the rest of the transverse colon, the descending colon, the sigmoid colon, and most of the rectum. Along the descending part of the duodenum, there is a potential watershed area between the celiac trunk blood supply and the superior mesenteric arterial blood supply. It is unusual for this area to become ischemic, whereas the watershed area between the superior mesenteric artery and the inferior mesenteric artery at the splenic flexure is extremely vulnerable to ischemia. In certain disease states, the region of the splenic flexure of the colon can become ischemic. When this occurs, the mucosa sloughs off, rendering the patient susceptible to infection and perforation of the large bowel, which then requires urgent surgical attention. Continues in the clinic Kant, figure 4.129. Arterial supply to the abdominal parts of the gastrointestinal system and to the spleen. In the clinic Kant, arteriosclerosis may occur throughout the abdominal aorta and at the openings of the celiac trunk and the superior mesenteric and inferior mesenteric arteries. Not infrequently, the inferior mesenteric artery becomes occluded. Interestingly, many of these patients do not suffer any complications because anastomosis between the right, middle, and left colic arteries gradually enlarge, forming a continuous marginal artery. The distal large bowel therefore becomes supplied by this enlarged marginal artery of Drummond, which replaces the blood supply of the inferior mesenteric artery, figure 4.130. If the openings of the celiac trunk and superior mesenteric artery become narrowed, the blood supply to the gut is diminished. After a heavy meal, the oxygen demand of the bowel therefore outstrips the limited supply of blood through the stenosed vessels, resulting in severe pain and discomfort, mesenteric angina. Patients with this condition tend not to eat because of the pain and rapidly lose weight. The diagnosis is determined by aortic angiography, and the stenoses of the celiac trunk and superior mesenteric artery are best appreciated in the lateral view. Fig. 4.130 enlarged marginal artery connecting the superior and inferior mesenteric arteries. Digital subtraction angiogram. Venous drainage. Venous drainage of the spleen, pancreas, gallbladder, and abdominal part of the gastrointestinal tract, except for the inferior part of the rectum, is through the portal system of veins, which deliver blood from these structures to the liver. Once blood passes through the hepatic sinusoids, it passes through progressively larger veins until it enters the hepatic veins, which return the venous blood to the inferior vena cava just inferior to the diaphragm. Portal vein. The portal vein is the final common pathway for transport of venous blood from the spleen, pancreas, gallbladder, and abdominal part of the gastrointestinal tract. It is formed by the union of the splenic vein and the superior mesenteric vein posterior to the neck of the pancreas at the level of vertebrae, figure 4.131. Ascending toward the liver, the portal vein passes posterior to the superior part of the duodenum and enters the right margin of the lesser omentum. As it passes through this part of the lesser omentum, it is anterior to the omental foramen and posterior to both the bile duct, which is slightly to its right, and the hepatic artery proper, which is slightly to its left. See figure 4.125 p347. On approaching the liver, the portal vein divides into right and left branches, which enter the liver parenchyma. Tributaries to the portal vein include and right and left gastric veins draining the lesser curvature of the stomach and abdominal esophagus, one cystic veins from the gallbladder, and the paraumbilical veins which are associated with the obliterated umbilical vein and connective veins on the anterior abdominal wall. Figure 4.133 on P357, splenic vein. The splenic vein forms from numerous smaller vessels, leaving the hilum of the spleen, figure 4.132. It passes to the right, passing through the splenorenal ligament with the splenic artery and the tail of the pancreas. Continuing to the right, the large straight splenic vein is in contact with the body of the pancreas as it crosses the posterior abdominal wall, posterior to the neck of the pancreas. The splenic vein joins the superior mesenteric vein to form the portal vein. Tributaries to the splenic vein include short gastric veins from the fundus and left part of the greater curvature of the stomach, paleptic at the left gastro-omental vein from the greater curvature of the stomach, in pancreatic veins draining the body and tail of the pancreas, and usually the inferior mesenteric vein, superior mesenteric vein. The superior mesenteric vein drains blood from the small intestine, cecum, ascending colon, and transverse colon, figure 4.132. It begins in the right iliac fossa as veins draining the terminal ileum, cecum, and appendix join, and ascends in the mesentery to the right of the superior mesenteric artery. Fig. 4.132 venous drainage of the abdominal portion of the gastrointestinal tract. Abdomen. Posterior to the neck of the pancreas, the superior mesenteric vein joins the splenic vein to form the portal vein, as a corresponding vein accompanies each branch of the superior mesenteric artery. Tributaries to the superior mesenteric vein include jejunal, ileal, ileocolic, right colic, and middle colic veins. Additional tributaries include the right gastro-omental vein, draining the right part of the greater curvature of the stomach, and the anterior and posterior inferior pancreatico-duodenal veins, which pass alongside the arteries of the same name. The anterior superior pancreatico-duodenal vein usually empties into the right gastro-omental vein, and the posterior superior pancreatico-duodenal vein usually empties directly into the portal vein. Inferior mesenteric vein. The inferior mesenteric vein drains blood from the rectum, sigmoid colon, descending colon, and splenic flexure, figure 4.132. It begins as the superior rectal vein in a sense, receiving tributaries from the sigmoid veins and the left colic vein. All these veins accompany arteries of the same name. Continuing to ascend, the inferior mesenteric vein passes posterior to the body of the pancreas and usually joins the splenic vein. Occasionally, it ends at the junction of the splenic and superior mesenteric veins, or joins the superior mesenteric vein. In the clinic, hepatic cirrhosis. Cirrhosis is a complex disorder of the liver, the diagnosis of which is confirmed histologically. When a diagnosis is suspected, a liver biopsy is necessary. Cirrhosis is characterized by widespread hepatic fibrosis, interspersed with areas of nodular regeneration and abnormal reconstruction of pre-existing lobular architecture. The presence of cirrhosis implies previous or continuing liver cell damage. The etiology of cirrhosis is complex and includes toxins, alcohol, viral inflammation, biliary obstruction, vascular outlet obstruction, nutritional malnutrition causes, and inherited anatomical and metabolic disorders. As the cirrhosis progresses, the intrahepatic vasculature is distorted, which in turn leads to increased pressure in the portal vein and its draining tributaries, portal hypertension. Portal hypertension produces increased pressure in the splenic venules, leading to splenic enlargement. At the sites of portosystemic anastomosis, see below, large dilated veins varices develop. These veins are susceptible to bleeding and may produce marked blood loss, which in some instances can be fatal. The liver is responsible for the production of numerous proteins, including those of the clotting cascade. Any disorder of the liver, including infection and cirrhosis, may decrease the production of these proteins and so prevent adequate blood clotting. Patients with severe cirrhosis of the liver have a significant risk of serious bleeding even from small cuts. In addition, when varices rupture, there is a danger of rapid exsanguination. As the liver progressively fails, the patient develops salt and water retention, which produces skin and subcutaneous edema. Fluid ascites is also retained in the peritoneal cavity, which can hold many liters. The poorly functioning liver cells, hepatocytes, are unable to break down blood and blood products, leading to an increase in the serum bilirubin level, which manifests as jaundice. With the failure of normal liver metabolism, toxic metabolic byproducts do not convert to non-toxic metabolites. This buildup of noxious compounds is made worse by the numerous portosystemic shunts, which allow the toxic metabolites to bypass the liver. Patients may develop severe neurological features called hepatic encephalopathy that can manifest as acute confusion, epileptic fits, or psychotic state. Hepatic encephalopathy is one of the urgent criteria for liver transplantation. If the condition is not reversed, it leads to irreversible neurological damage and death. Portosystemic anastomosis. The hepatic portal system drains blood from the visceral organs of the abdomen to the liver. In normal individuals, 100% of the portal venous blood flow can be recovered from the hepatic veins, whereas in patients with elevated portal vein pressure, e.g. from cirrhosis, there is significantly less blood flow to the liver. The rest of in the clinic can't. Blood enters collateral channels, which drain into the systemic circulation at specific points. Figure 41133. The largest of these collaterals occur at the gastroesophageal junction around the cardia of the stomach, where the left gastric vein and its tributaries form a portosystemic anastomosis with tributaries to the azygos system of veins of the caval system, and the anus, the superior rectal vein of the portal system, anastomoses with the middle and inferior rectal veins of the systemic venous system, and the anterior abdominal wall around the umbilicus, the para-umbilical veins anastomose with veins on the anterior abdominal wall. When the pressure in the portal vein is elevated, venous enlargement varices tend to occur at and around the sites of portosystemic anastomoses, and these enlarged veins are called varices at the anorectal junction, esophageal varices at the gastroesophageal junction, and caput medusae at the umbilicus. Esophageal varices are susceptible to trauma and, once damaged, may bleed profusely, requiring urgent surgical intervention. Fig. 4.133 Portosystemic anastomosis. Lymphatics. Lymphatic drainage of the abdominal part of the gastrointestinal tract, as low as the inferior part of the rectum, as well as the spleen, pancreas, gallbladder, and liver, is through vessels and nodes that eventually end in large collections of pre-aortic lymph nodes at the origins of the three anterior branches of the abdominal aorta, which supply these structures. These collections are therefore referred to as the celiac, superior mesenteric, and inferior mesenteric groups of pre-aortic lymph nodes. Lymph from viscera is supplied by three routes: the celiac trunk, i.e. structures that are part of the abdominal foregut, drains to pre-aortic nodes near the origin of the celiac trunk, figure 4.134. These celiac nodes also receive lymph from the superior mesenteric and inferior mesenteric groups of pre-aortic nodes, and lymph from the celiac nodes enters the cisterna chyli, the superior mesenteric artery, i.e. structures that are part of the abdominal midgut, drains to pre-aortic nodes near the origin of the superior mesenteric artery, fig. 134. These superior mesenteric nodes also receive lymph from the inferior mesenteric groups of pre-aortic nodes, and lymph from the superior mesenteric nodes drains to the celiac nodes, the inferior mesenteric artery, i.e. structures that are part of the abdominal hindgut, drains to pre-aortic nodes near the origin of the inferior mesenteric artery, figure 4.134, and lymph from the inferior mesenteric nodes drains to the superior mesenteric nodes. Innervation. Abdominal viscera are innervated by both extrinsic and intrinsic components of the nervous system. Intrinsic innervation involves receiving motor impulses from and sending sensory information to the central nervous system. Intrinsic innervation involves the regulation of digestive tract activities by a generally self-sufficient network of sensory and motor neurons, the enteric nervous system. Abdominal viscera receiving extrinsic innervation include the abdominal part of the gastrointestinal tract, the spleen, the pancreas, the gallbladder, and the liver. These viscera send sensory information back to the central nervous system through visceral afferent fibers and receive motor impulses from the central nervous system through visceral efferent fibers. Fig. 4.134. Lymphatic drainage of the abdominal portion of the gastrointestinal tract. The visceral efferent fibers are part of the sympathetic and parasympathetic parts of the autonomic division of the peripheral nervous system. Structural components serving as conduits for these afferent and efferent fibers include posterior and anterior roots of the spinal cord, respectively, spinal nerves, anterior rami, white and gray rami communicantes, the sympathetic trunks, splanchnic nerves carrying sympathetic fibers, thoracic, lumbar, and sacral, parasympathetic fibers, pelvic, the prevertebral plexus and related ganglia, and the vagus nerves X. The enteric nervous system consists of motor and sensory neurons in two interconnected plexuses in the walls of the gastrointestinal tract. These neurons control the coordinated contraction and relaxation of intestinal smooth muscle and regulate gastric secretion and blood flow. Sympathetic trunks. The sympathetic trunks are two parallel nerve cords extending on either side of the vertebral column from the base of the skull to the coccyx, figure 4.135. As they pass through the neck, they lie posterior to the carotid sheath. In the upper thorax, they are anterior to the necks of the ribs, while in the lower thorax they are on the lateral. Fig. 4.135 Sympathetic trunks. Aspect of the vertebral bodies. In the abdomen, they are anterolateral to the lumbar vertebral bodies, and continuing into the pelvis, they are anterior to the sacrum. The two sympathetic trunks come together anterior to the coccyx to form the ganglion impar. Throughout the extent of the sympathetic trunks, small raised areas are visible. These collections of neuronal cell bodies outside the CNS are the paravertebral sympathetic ganglia. There are usually 3 ganglia in the cervical region and 11 or 12 ganglia in the thoracic region, station 4 ganglia in the lumbar region, ganglia in the sacral region, 4 or 5 ganglia in the sacral region, and ganglion impar anterior to the coccyx, figure 4.135. The ganglia and trunks are connected to adjacent spinal nerves by gray rami communicantes throughout the length of the sympathetic trunk and by white rami communicantes in the thoracic and upper lumbar parts of the trunk 1 to L2. Neuronal fibers found in the sympathetic trunks include preganglionic and postganglionic sympathetic fibers and visceral afferent fibers. Splanchnic nerves. The splanchnic nerves are important components in the innervation of the abdominal viscera. They pass from the sympathetic trunk or sympathetic ganglia associated with the trunk to the prevertebral plexus and ganglia anterior to the abdominal aorta. There are 2 different types of splanchnic nerves depending on the type of visceral efferent fiber they are carrying. The thoracic, lumbar, and sacral splanchnic nerves carry preganglionic sympathetic fibers from the sympathetic trunk to ganglia in the prevertebral plexus and also visceral afferent fibers. The pelvic splanchnic nerves carry preganglionic parasympathetic fibers from anterior rami of S2, S3, and S. Spinal nerves to an extension of the prevertebral plexus in the pelvis. The inferior hypogastric plexus or pelvic plexus. Thoracic splanchnic nerves. 3 thoracic splanchnic nerves pass from sympathetic ganglia along the sympathetic trunk in the thorax to the prevertebral plexus and ganglia associated with the abdominal aorta. Abdomen figure 44136. The greater splenic nerve arises from the 5th to the 9th or 10th thoracic ganglia and travels to the celiac ganglion in the abdomen, a prevertebral ganglion associated with the celiac trunk. The lesser splenic nerve arises from the 9th and 10th or 10th and 11th thoracic ganglia and travels to the aortic-renal ganglion, and the least splenic nerve, when present, arises from the 12th thoracic ganglion and travels to the renal plexus. Lumbar and sacral splenic nerves. There are usually 2 to 4 lumbar splenic nerves, which pass from the lumbar part of the sympathetic trunk or associated ganglia and enter the prevertebral plexus, figure 4.136. Similarly, the sacral splenic nerves pass from the sacral part of the sympathetic trunk or associated ganglia and enter the inferior hypogastric plexus, which is an extension of the prevertebral plexus, into the pelvis. Pelvic splenic nerves. The pelvic splenic nerves, parasympathetic root, are unique. They are the only splenic nerves that carry parasympathetic fibers. In other words, they do not originate from the sympathetic trunks. Rather, they originate directly from the anterior rami of S2 to S4. Preganglionic parasympathetic fibers originating in the sacral spinal cord pass from the S2 to S4 spinal nerves to the inferior hypogastric plexus, figure 4.136. Once in this plexus, some of these fibers pass upward, enter the abdominal prevertebral plexus, and distribute with the arteries supplying the hindgut. This provides the pathway for innervation of the distal 1/3 of the transverse colon, the descending colon, and the sigmoid colon by preganglionic parasympathetic fibers, abdominal prevertebral plexus, and ganglia. The abdominal prevertebral plexus is a collection of nerve fibers that surrounds the abdominal aorta and is continuous onto its major branches. Scattered throughout the length of the abdominal prevertebral plexus are cell bodies of postganglionic sympathetic fibers. Some of these cell bodies are organized into distinct ganglia, while others are more random in their distribution. The ganglia are usually associated with specific branches of the abdominal aorta and named after these branches. The 3 major divisions of the abdominal prevertebral plexus and associated ganglia are the celiac, aortic, and superior hypogastric plexuses, figure 4.137. The celiac plexus is the large accumulation of nerve fibers and ganglia associated with the roots of the celiac trunk and superior mesenteric artery immediately below the aortic hiatus of the diaphragm. Ganglia associated with the celiac plexus include 2 celiac ganglia, a single superior mesenteric ganglion, and 2 aortic-renal ganglia. The aortic plexus consists of nerve fibers and associated ganglia on the anterior and lateral surfaces of the abdominal aorta, extending from just below the origin of the superior mesenteric artery to the bifurcation of the aorta into the 2 common iliac arteries. The major ganglion in this plexus is the inferior mesenteric ganglion at the root of the inferior mesenteric artery. The superior hypogastric plexus contains numerous small ganglia and is the final part of the abdominal prevertebral plexus before the prevertebral plexus continues into the pelvic cavity. Each of these major plexuses gives origin to a number of secondary plexuses, which may also contain small ganglia. These plexuses are usually named after the vessels with which they are associated. For example, the celiac plexus is usually described as giving origin to the superior mesenteric plexus and the renal plexus, as well as other plexuses that extend out along the various branches of the celiac trunk. Similarly, the aortic plexus has secondary plexuses consisting of the inferior mesenteric plexus, the spermatic plexus, and the external iliac plexus. Inferiorly, the superior hypogastric plexus divides into the hypogastric nerves, which descend into the pelvis and contribute to the formation of the inferior hypogastric or pelvic plexus, figure 4.137. The abdominal prevertebral plexus receives and preganglionic, parasympathetic, and visceral afferent fibers from the vagus nerves, X, and preganglionic, sympathetic, and visceral afferent fibers from the thoracic and lumbar splanchnic nerves, and preganglionic, parasympathetic fibers from the pelvic splanchnic nerves. Parasympathetic innervation. Parasympathetic innervation of the abdominal part of the gastrointestinal tract and of the spleen, pancreas, gallbladder, and liver is from two sources: the vagus nerves X and the pelvic splanchnic nerves. Fig. 4.137. Abdominal prevertebral plexus and ganglia. Vagus nerves. The vagus nerves X enter the abdomen associated with the esophagus. As the esophagus passes through the diaphragm, figure 4.138, and provide parasympathetic innervation to the foregut and midgut. After entering the abdomen as the anterior and posterior vagal trunks, they send branches to the abdominal prevertebral plexus. These branches contain preganglionic parasympathetic fibers and visceral afferent fibers, which are distributed with the other components of the prevertebral plexus along the branches of the abdominal aorta. Pelvic splanchnic nerves. The pelvic splanchnic nerves, carrying preganglionic parasympathetic fibers from S2 to S4 spinal cord levels, enter the inferior hypogastric plexus in the pelvis. Some of these fibers move upward into the inferior mesenteric part of the prevertebral plexus in the abdomen, figure 4.138. Once there, these fibers are distributed with branches of Fig. 4.138, parasympathetic innervation of the abdominal portion of the gastrointestinal tract, the inferior mesenteric artery, and provide parasympathetic innervation to the hindgut. Enteric system. The enteric system is a division of the visceral part of the nervous system and is a local neuronal circuit in the wall of the gastrointestinal tract. It consists of motor and sensory neurons organized into two interconnected plexuses. The myenteric and submucosal plexus is between the layers of the gastrointestinal wall, and the associated nerve fibers that pass between the plexuses and from the plexuses to the adjacent tissue, figure 4.139. The enteric system regulates and coordinates numerous gastrointestinal tract activities, including gastric secretory activity, gastrointestinal blood flow, and the contraction and relaxation cycles of smooth muscle peristalsis. Although the enteric system is generally independent of the central nervous system, it does receive input from postganglionic sympathetic and preganglionic parasympathetic neurons that modifies its activities. Sympathetic innervation of the stomach. The pathway of sympathetic innervation of the stomach is as follows. A preganglionic sympathetic fiber originating at the T6 level of the spinal cord enters an anterior route to leave the spinal cord. At the level of the intervertebral foramen, the anterior root, which contains the preganglionic fiber, and a posterior root join to form a spinal nerve. Outside the vertebral column, the preganglionic fiber leaves the anterior ramus of the spinal nerve through the white ramus communicans. The white ramus communicans, containing the preganglionic fiber, connects to the sympathetic trunk. Entering the sympathetic trunk, the preganglionic fiber does not synapse but passes through the trunk and enters the greater splanchnic nerve. The greater splanchnic nerve passes through the crura of the diaphragm and enters the celiac ganglion. In the celiac ganglion, the preganglionic fiber synapses with the postganglionic neuron. The postganglionic fiber joins the plexus of nerve fibers surrounding the celiac trunk and continues along its branches. The postganglionic fiber travels through the plexus of nerves accompanying the branches of the celiac trunk supplying the stomach and eventually reaches its point of distribution. This input from the sympathetic system may modify the activities of the gastrointestinal tract controlled by the enteric nervous system. In the clinic, surgery for obesity. Surgery for obesity is also known as weight loss surgery and bariatric surgery. This type of surgery has become increasingly popular over the last few years. For patients who are unable to achieve significant weight loss, through appropriate diet modification and exercise programs. It is often regarded as a last resort. Importantly, we have to recognize the increasing medical impact that overweight patients pose. With obesity, the patient is more likely to develop diabetes and cardiovascular problems and may suffer from increased general health disorders. All of these have a significant impact on healthcare budgeting and are regarded as serious conditions for the health of a nation. There are a number of surgical options to treat obesity. Surgery for patients who are morbidly obese can be categorized into two main groups: malabsorptive procedures and restrictive procedures. Malabsorptive procedures. There are a variety of bypass procedures that produce a malabsorption state, preventing further weight gain and also producing weight loss. There are complications which may include anemia, osteoporosis, and diarrhea, e.g. jejunum bypass. Predominantly restrictive procedures. Restrictive procedures involve placing a band or stapling in or around the stomach to decrease the size of the organ. This reduction produces an earlier feeling of satiety and prevents the patient from overeating. Combination procedure. Probably the most popular procedure currently in the United States is gastric bypass surgery. This procedure involves stapling the proximal stomach and joining a loop of small bowel to the small gastric remnant. The procedure is usually performed by fashioning a Roux-en-Y loop with alimentary and pancreatico-biliary limbs. The other type of the procedure, sleeve gastrectomy, is increasing in popularity because it can be used in patients deemed to be at high risk for gastric bypass surgery. It involves reduction of the gastric lumen by removing a large portion of the stomach along the greater curvature. Any overweight patient undergoing surgery faces significant risk and increased morbidity, with mortality rates from 1% to 5%. Posterior abdominal region. The posterior abdominal region is posterior to the abdominal part of the gastrointestinal tract, the spleen, and the pancreas, figure 4.140. This area, bounded by bones and muscles making up the posterior abdominal wall, contains numerous structures that not only are directly involved in the activities of the abdominal contents, but also use this area as a conduit between body regions. Examples include the abdominal aorta and its associated nerve plexuses, the inferior vena cava, the sympathetic trunks, and lymphatics. There are also structures originating in this area that are critical to the normal function of other regions of the body, i.e., the lumbar plexus of nerves, and there are organs that associate with this area during development and remain in it in the adult, i.e., the kidneys and suprarenal glands. Posterior abdominal wall bones, lumbar vertebrae, and the sacrum. Projecting into the midline of the posterior abdominal area are the bodies of the 5 lumbar vertebrae. Figure 4.141. The prominence of these structures in this region is due to the secondary curvature, a forward convexity of the lumbar part of the vertebral column. The lumbar vertebrae can be distinguished from cervical and thoracic vertebrae because of their size. They are much larger than any other vertebrae in any other region. The vertebral bodies are massive and progressively increase in size from vertebrae to LV. The pedicles are short and stocky. The transverse processes are long and slender, and the spinous processes are large and stubby. The articular processes are large and oriented medially and laterally, which promotes flexion and extension in this part of the vertebral column. Between each lumbar vertebra is an intervertebral disc, which completes this part of the midline boundary of the posterior abdominal wall. The midline boundary of the posterior abdominal wall, inferior to the lumbar vertebrae, consists of the upper margin of the sacrum, figure 4.141. The sacrum is formed by the fusion of the 5 sacral vertebrae into a single wedge-shaped bony structure that is broad superiorly and narrows inferiorly. Its concave anterior surface and its convex posterior surface contain anterior and posterior sacroforamina for the anterior and posterior rami of spinal nerves to pass through. Pelvic bones. The ilia, which are components of each pelvic bone, attach laterally to the sacrum at the sacroiliac joints, figure 4.141. The upper part of each ilium expands outward into a thin wing-like area, the iliac fossa. The medial side of this region of each iliac bone and the related muscles are components of the posterior abdominal wall. Ribs, superiorly ribs G and Chua, complete the bony framework of the posterior abdominal wall, Fig 4. These ribs are unique in that they do not articulate with the sternum or other ribs. They have a single articular facet on their heads, and they do not have necks or tubercles. Rib G is posterior to the superior part of the left kidney, and rib swell is posterior to the superior part of both kidneys. Also, rib swell serves as a point of attachment for numerous muscles and ligaments. Abdomen muscles. Muscles forming the medial, lateral, inferior, and superior boundaries of the posterior abdominal region fill in the bony framework of the posterior abdominal wall, Table 4.2. Medially are the psoas major and minor muscles. Laterally is the quadratus lumborum muscle. Inferiorly is the iliacus muscle, and superiorly is the diaphragm, Figs. 4.142 and 4.143. Psoas major and minor. Medially, the psoas major muscles cover the anterolateral surface of the bodies of the lumbar vertebrae, filling in the space between the vertebral bodies and the transverse processes, Figure 4.142. Each of these muscles arises from the bodies of vertebra TXI and all 5 lumbar vertebrae, from the intervertebral discs between each vertebra, and from the transverse processes of the lumbar vertebrae. Passing inferiorly along the pelvic brim, each muscle continues into the anterior thigh under the inguinal ligament to attach to the lesser trochanter of the femur. The psoas major muscle flexes the thigh at the hip joint when the trunk is stabilized, and flexes the trunk against gravity when the body is supine. It is innervated by anterior rami of nerves L1 to L3. Associated with the psoas major muscle is the psoas minor muscle, which is sometimes absent. Lying on the surface of the psoas major when present, this slender muscle arises from vertebrae texani and the intervening intervertebral disc. Its long tendon inserts into the pectinal line of the pelvic brim and the iliopubic eminence. Table 4.2. Muscle psoas major, psoas minor, quadratus lumborum, iliacus, posterior abdominal wall, muscles origin, lateral surface of bodies of TXII, and lead to LV vertebrae, transverse processes of the lumbar vertebrae, and the intervertebral discs between TXII and lead to LV vertebrae. Lateral surface of bodies of TXII and lead vertebrae, an intervening intervertebral disc transverse process of LV vertebra, iliolumbar ligament, and iliac. Crest upper 2/3 of iliac fossa, anterior sacroiliac and iliolumbar ligaments, and upper lateral surface of sacrum insertion, lesser trochanter of the femur, pectineal line of the pelvic brim, and iliopubic eminence transverse processes of lead to live vertebrae and inferior border of rib swell, lesser trochanter of femur innervation, anterior rami of L1 to L3, anterior rami of L1, anterior rami of D12, and L1 to L4. Femoral nerve, L2 to L4, function flexion of thigh at hip joint, weak flexion of lumbar vertebral column depress, and stabilize rib swell, and some lateral bending of trunk flexion of thigh at hip joint. The psoas minor is a weak flexor of the lumbar vertebral column and is innervated by the anterior ramus of nerve L1, quadratus lumborum. Laterally, the quadratus lumborum muscles fill the space between rib swell and the iliac crest on both sides of the vertebral column, Figure 4.142. They are overlapped medially by the psoas major muscles. Along their lateral borders are the transversus abdominis muscles. Each quadratus lumborum muscle arises from the transverse process of vertebra LV, the iliolumbar ligament, and the adjoining part of the iliac crest. The muscle attaches superiorly to the transverse process of the first 4 lumbar vertebrae and the inferior border of rib. 12th, the quadratus lumborum muscles depress and stabilize the 12th ribs and contribute to lateral bending of the trunk. Acting together, the muscles may extend the lumbar part of the vertebral column. They are innervated by anterior rami of T12 and L1 to L4 spinal nerves, iliacus. Inferiorly, an iliacus muscle fills the iliac fossa on each side, figure 4.142. From this expansive origin covering the iliac fossa, the muscle passes inferiorly, joins with the psoas major muscle, and attaches to the lesser trochanter of the femur. As they pass into the thigh, these combined muscles are referred to as the iliopsoas muscle. Like the psoas major muscle, the iliacus flexes the thigh, the hip joint, when the trunk is stabilized, and flexes the trunk against gravity when the body is supine. It is innervated by branches of the femoral nerve, diaphragm. Superiorly, the diaphragm forms the boundary of the posterior abdominal region. This musculotendinous sheet also separates the abdominal cavity from the thoracic cavity. Structurally, the diaphragm consists of a central tendinous part into which the circumferentially arranged muscle fibers attach, figure 4.143. The diaphragm is abdomen. Anchored to the lumbar vertebrae by musculotendinous crura, which blend with the anterior longitudinal ligament of the vertebral column, the right crus is the longest and broadest of the crura and is attached to the bodies of vertebrae li to li and the intervening intervertebral discs, figure 4.144. Similarly, the left crus is attached to vertebrae li and lii and the associated intervertebral disc. The crura are connected across the midline by a tendinous arch, the median arcuate ligament, which passes anterior to the aorta, figure 4.144. Lateral to the crura, a second tendinous arch is formed by the fascia covering the upper part of the psoas major muscle. This is the medial arcuate ligament, which is attached medially to the sides of vertebrae li and laterally to the transverse process of vertebra li, figure 4.144. A third tendinous arch, the lateral arcuate ligament, is formed by a thickening in the fascia that covers the quadratus lumborum. It is attached medially to the transverse process of vertebra li and laterally to rib south, figure 4.144. The medial and lateral arcuate ligaments serve as points of origin for some of the muscular components of the diaphragm, structures passing through or around the diaphragm. Numerous structures pass through or around the diaphragm, figure 4.143. The aorta passes posterior to the diaphragm and anterior to the vertebral bodies. At the lower level of vertebra TXI, it is between the two crura of the diaphragm and posterior to the median arcuate ligament, just to the left of midline. Accompanying the aorta through the aortic hiatus is the thoracic duct and sometimes the azygos vein. The esophagus passes through the musculature of the right crus of the diaphragm at the level of vertebra TX, just to the left of the aortic hiatus. Passing through the esophageal hiatus with the esophagus of the interior and posterior vagal trunks, the esophageal branches of the left gastric artery and vein, and a few lymphatic vessels. And the third large opening in the diaphragm is the caval opening, through which the inferior vena cava passes from the abdominal cavity to the thoracic cavity, figure 4.143 at approximately vertebra TVI, in the central tendinous part of the diaphragm. Accompanying the inferior vena cava through the caval opening is the right phrenic nerve. The left phrenic nerve passes through the muscular part of the diaphragm just anterior to the central tendon on the left side. Additional structures pass through small openings either in or just outside the diaphragm as they pass from the thoracic cavity to the abdominal cavity. Figure 4. The greater, lesser, and least, when present, splanchnic nerves pass through the crura on either side. The hemiazygos vein passes through the left crus, and passing posterior to the medial arcuate ligament on either side are the sympathetic trunks. In passing anterior to the diaphragm, just deep to the ribs, are the superior epigastric vessels. And other vessels and nerves i.e., the musculophrenic vessels and intercostal nerves, also pass through the diaphragm at various points. Domes, the classic appearance of the right and left domes of the diaphragm, is caused by the underlying abdominal contents pushing these lateral areas upward and by the fibrous pericardium, which is attached centrally, causing a flattening of the diaphragm. In this area, figure 4.145, the domes are produced by the liver on the right, with some contribution from the right kidney and the right suprarenal gland, and the fundus of the stomach and spleen on the left, with contributions from the left kidney and the left suprarenal gland. Although the height of these domes varies during breathing, a reasonable estimate in normal expiration places the left dome at the fifth intercostal space and the right dome at rib fifth. This is important to remember when percussing the thorax. During inspiration, the muscular part of the diaphragm contracts, causing the central tendon of the diaphragm to be drawn inferiorly. This results in some flattening of the figure 4.145 right and left domes of the diaphragm. Chest radiograph. Domes, enlargement of the thoracic cavity, and a reduction in intrathoracic pressure. The physiological effect of these changes is that air enters the lungs and venous return to the heart is enhanced. Blood supply. There is blood supply to the diaphragm on its superior and inferior surfaces. Superiorly, the musculophrenic and pericardiophrenic arteries, both branches of the internal thoracic artery, and the superior phrenic artery, a branch of the thoracic aorta, supply the diaphragm. Inferiorly, the inferior phrenic arteries, branches of the abdominal aorta, supply the diaphragm. See figure 4.143. Venous drainage is through companion veins to these arteries. Innervation. Innervation of the diaphragm is primarily by the phrenic nerves. These nerves, from the C3 to C5 spinal cord levels, provide all motor innervation to the diaphragm and sensory fibers to the central part. They pass through the thoracic cavity between the mediastinal pleura and the pericardium to the superior surface of the diaphragm. At this point, the right phrenic nerve accompanies the inferior vena cava through the diaphragm, and the left phrenic nerve passes through the diaphragm by itself. See figure 4.143. Additional sensory fibers are supplied to the peripheral areas of the diaphragm by intercostal nerves. In the clinic, psoas muscle abscess, at first glance, it is difficult to appreciate why the psoas muscle sheath is of greater importance than any other muscle sheath. The psoas muscle and its sheath arise not only from the lumbar vertebrae, but also from the intervertebral discs between each vertebra. This disc origin is of critical importance. In certain types of infection, the intervertebral disc is preferentially affected, e.g. tuberculosis and salmonella discitis. As the infection of the disc develops, the infection spreads anteriorly and anterolaterally. In the anterolateral position, the infection passes into psoas muscle sheath and spreads within the muscle and sheath and may appear below the inguinal ligament as a mass. In the clinic, diaphragmatic hernias. To understand why a hernia occurs through the diaphragm, it is necessary to consider the embryology of the diaphragm. The diaphragm is formed from four structures: the septum transversum, the posterior esophageal mesentery, the pleuroperitoneal membrane, and the peripheral rim, which eventually fuse together, separating the abdominal cavity from the thoracic cavity. The septum transversum forms the central tendon, which develops from a mesodermal origin superior to the embryo's head, and then moves to its more adult position during folding of the cephalic portion of the embryo. Fusion of the various components of the diaphragm may fail, and hernias may occur through the failed points of fusion. Figure 4.146. The commonest sites are between the xiphoid process and the costal margins on the right, Morgani's hernia, and through an opening on the left when the pleuroperitoneal membrane fails to close the pericardioperitoneal canal, Bochdolek's hernia. Hernias may also occur through the central tendon, and through a congenitally large esophageal hiatus. Morgagni's and Bogdalik's hernias tend to appear at or around the time of birth or in early infancy. They allow abdominal bowel to enter the thoracic cavity, which may compress the lungs and reduce respiratory function. Most of these hernias require surgical closure of the diaphragmatic defect. However, large hernias can lead to pulmonary hypoplasia, and the long-term outcome depends more on the degree of the hypoplasia rather than on the surgical repair itself. Occasionally, small defects within the diaphragm fail to permit bowel through, but do allow free movement of fluid. Patients with ascites may develop pleural effusions, while patients with pleural effusions may develop ascites when these defects are present. In the clinic, hiatal hernia. At the level of the esophageal hiatus, the diaphragm may be lax, allowing the fundus of the stomach to herniate into the posterior mediastinum in 4.148. This typically causes symptoms of acid reflux. Ulceration may occur and may produce bleeding and anemia. The diagnosis is usually made by barium studies or endoscopy. Hiatal hernia is often asymptomatic and is frequently found incidentally on CT imaging performed for unrelated complaints. Treatment in the first instance is by medical management, although surgery may be necessary. Gastroesophageal junction. Figure 4.147, lower esophagus and upper stomach showing a hiatal hernia. Radiograph using barium. Figure 4.148, coronal CT of hiatal hernia. Viscera. Kidneys. The bean-shaped kidneys are retroperitoneal in the posterior abdominal region, figure 4.149. They lie in the extraperitoneal connective tissue immediately lateral to the vertebral column. In the supine position, the kidneys extend from approximately vertebra texii superiorly to vertebra alae inferiorly, with the right kidney somewhat lower than the left because of its relationship with the liver. Although they are similar in size and shape, the left kidney is a longer and more slender organ than the right kidney and nearer to the midline. Relationships to other structures. The anterior surface of the right kidney is related to numerous structures, some of which are separated from the kidney by a layer of peritoneum, and some of which are directly against the kidney, figure 4.150. A small part of the superior pole is covered by the right suprarenal gland, and moving inferiorly, a large part of the rest of the upper part of the anterior surface is against the liver and is separated from it by a layer of peritoneum. Medially, the descending part of the duodenum is retroperitoneal and contacts the kidney. The inferior pole of the kidney on its lateral side is directly associated with the right colic flexure and, on its medial side, is covered by a segment of the intraperitoneal small intestine. The anterior surface of the left kidney is also related to numerous structures, some with an intervening layer of peritoneum and some directly against the kidney, figure 4.150. A small part of the superior pole on its medial side is covered by the left suprarenal gland, and the rest of the superior pole is covered by the intraperitoneal stomach and spleen. When moving inferiorly, the retroperitoneal pancreas covers the middle part of the kidney. On its lateral side, the lower half of the kidney is covered by the left colic flexure and the beginning of the descending colon, and on its medial side, by the parts of the intraperitoneal jejunum. Posteriorly, the right and left kidneys are related to similar structures, figure 4.151. Superiorly is the diaphragm, and inferior to this, moving in a medial to lateral direction, are the psoas major, quadratus lumborum, and transversus abdominis muscles. The superior pole of the right kidney is anterior to ribs well, while the same region of the left kidney is anterior to ribs she and 12th pleural sacs, and specifically the costodiaphragmatic recesses therefore extend posterior to the kidneys. Also passing posterior to the kidneys are the subcostal vessels and nerves, and the iliohypogastric and ilioinguinal nerves, renal fat and fascia. The kidneys are enclosed in and associated with a unique arrangement of fascia and fat. Immediately outside the renal capsule, there is an accumulation of extraperitoneal fat, the perinephric fat, perirenal fat, which completely surrounds the kidney, figure 4.152. Enclosing the perinephric fat is a membranous condensation of the extraperitoneal fascia, the renal fascia. The suprarenal glands are also enclosed in this fascial compartment, usually separated from the kidneys by a thin septum. The renal fascia must be incised in any surgical approach to this organ. At the lateral margins of each kidney, the anterior and posterior layers of the renal fascia fuse, figure 4.152. This fused layer may connect with the transversalis fascia on the lateral abdominal wall. Above each suprarenal gland, the anterior and posterior layers of the renal fascia fuse and blend with the fascia that covers the diaphragm. Medially, the anterior layer of the renal fascia continues over the vessels in the hilum and fuses with the connective tissue associated with the abdominal aorta and the inferior vena cava, figure 4.152. In some cases, the anterior layer may cross the midline to the opposite side and blend with its companion layer. The posterior layer of the renal fascia passes medially between the kidney and the fascia covering the quadratus lumborum muscle to fuse with the fascia covering the psoas major muscle. Inferiorly, the anterior and posterior layers of the renal fascia enclose the ureters. In addition to perinephric fat in the renal fascia, a final layer of perinephric fat, perirenal fat, completes the fat and fascias associated with the kidney, figure 4.152. This fat accumulates posterior and posterolateral to each kidney. Figure 4.152 organization of fat and fascia surrounding the kidney. Kidney structure. Each kidney has a smooth anterior and posterior surface covered by a fibrous capsule, which is easily removable except during disease. On the medial margin of each kidney is the hilum of the kidney, which is a deep vertical slit through which renal vessels, lymphatics, and nerves enter and leave the substance of the kidney, figure 4.153. Internally, the hilum is continuous with the renal sinus. Perinephric fat continues into the hilum and sinus and surrounds all structures. Each kidney consists of an outer renal cortex and an inner renal medulla. The renal cortex is a continuous band of pale tissue that completely surrounds the renal medulla. Extensions of the renal cortex, the renal columns project, into the inner aspect of the kidney, dividing the renal medulla into discontinuous aggregations of triangular-shaped tissue, the renal pyramids. The bases of the renal pyramids are directed outward toward the renal cortex, while the apex of each renal pyramid projects inward toward the renal sinus. The apical projection renal papilla contains the openings of the papillary ducts draining the renal tubules and is surrounded by a minor calyx. The minor calyces receive urine from the papillary ducts and represent the proximal parts of the tube that will eventually form the ureter, figure 4.153. In the renal sinus, several minor calyces unite to form a major calyx, and 2 or 3 major calyces unite to form the renal pelvis, which is the funnel-shaped superior end of the ureters, renal vasculature, and lymphatics. A single large renal artery, a lateral branch of the abdominal aorta, supplies each kidney. These vessels usually arise just inferior to the origin of the superior mesenteric artery between vertebrae and Lee, figure 4.154. The left renal artery usually arises a little higher than the right, and the right renal artery is longer and passes posterior to the inferior vena cava. As each renal artery approaches the renal hilum, it divides into anterior and posterior branches which supply the renal parenchyma. Accessory renal arteries are common. They originate from the lateral aspect of the abdominal aorta, either above or below the primary renal arteries, enter the hilum with the primary arteries, or pass directly into the kidney at some other level, and are commonly called extrahilar arteries. Multiple renal veins contribute to the formation of the left and right renal veins, both of which are anterior to the renal arteries, figure 4.154a. Importantly, the longer left renal vein crosses the midline anterior to the abdomen. aorta, and posterior to the superior mesenteric artery, and can be compressed by an aneurysm in either of these two vessels, figure 4.154b. The lymphatic drainage of each kidney is to the lateral aortic lumbar nodes around the origin of the renal artery. Ureters. The ureters are muscular tubes that transport urine from the kidneys to the bladder. They are continuous superiorly with the renal pelvis, which is a funnel-shaped structure in the renal sinus. The renal pelvis is formed from a condensation of 2 or 3 major calyces, which in turn are formed by the condensation of several minor calyces, see figure 4.153. The minor calyces surround a renal papilla. The renal pelvis narrows as it passes inferiorly through the hilum of the kidney and becomes continuous with the ureter at the uretero-pelvic junction, figure 4.155. Inferior to this junction, the ureters descend retroperitoneally on the medial aspect of the psoas major muscle. At the pelvic brim, the ureters cross either the end of the common iliac artery or the beginning of the external iliac artery, enter the pelvic cavity, and continue their journey to the bladder. At 3 points along their course, the ureters are constricted, figure 4.155. The first point is at the uretero-pelvic junction. The second point is where the ureters cross the common iliac vessels at the pelvic brim. The third point is where the ureters enter the wall of the bladder. Kidney stones can become lodged at these constrictions. Ureteric vasculature and lymphatics. The ureters receive arterial branches from adjacent vessels as they pass toward the bladder, figure 4.155. The renal arteries supply the upper end. The middle part may receive branches from the abdominal aorta, the testicular or ovarian arteries, and the common iliac arteries. In the pelvic cavity, the ureters are supplied by one or more arteries from branches of the internal iliac arteries. In all cases, arteries reaching the ureters divide into ascending and descending branches, which form longitudinal anastomoses. In the clinic, urinary tract stones calculi occur more frequently in men than in women, are most common in people aged between 20 and 60 years, and are usually associated with sedentary lifestyles. The stones are polycrystalline aggregates of calcium, phosphate, oxalate, urate, and other soluble salts within an organic matrix. The urine becomes saturated with these salts, and small variations in the pH cause the salts to precipitate. Typically, the patient has pain that radiates from the infrascapular region, low and into the groin, and even into the scrotum or labia majora. Blood in the urine hematuria may also be noticed. Infection must be excluded because certain species of bacteria are commonly associated with urinary tract stones. The complications of urinary tract stones include infection, urinary obstruction, and renal failure. Stones may also develop within the bladder and produce marked irritation, causing pain and discomfort. The diagnosis of urinary tract stones is based upon history and examination. Stones are often visible on abdominal radiographs. Special investigations include ultrasound scanning, which may demonstrate the dilated renal pelvis and calyces when the urinary system is obstructed. This is the preferred way of imaging in pregnant women or when clinical suspicion is low. Low-dose CT of the urinary tract, CT cup, which allows the detection of even smaller stones, shows the exact level of obstruction and based on the size, density, and lymphatic drainage of the ureters follows a pattern similar to that of the arterial supply. Lymph from the upper part of each ureter drains to the lateral aortic lumbar nodes. The middle part of each ureter drains to lymph nodes associated with the common iliac vessels, and the inferior part of each ureter drains to lymph nodes associated with the external and internal iliac vessels. Ureteric innervation. Ureteric innervation is from the renal, aortic, superior hypogastric, and inferior hypogastric plexuses through nerves that follow the blood vessels. Visceral efferent fibers come from both sympathetic and parasympathetic sources. whereas visceral afferent fibers return to T11 to L2 spinal cord levels. Ureteric pain, which is usually related to distension of the ureter, is therefore referred to cutaneous areas supplied by T11 to L2 spinal cord levels. These areas would most likely include the posterior and lateral abdominal wall below the ribs and above the iliac crest, the pubic region, the scrotum in males, the labia majora in females, and the proximal anterior aspect of the thigh. Location of the stone can help the urologist plan a procedure to remove the stone. If necessary, extracorporeal shockwave lithotripsy versus ureteroscopy, percutaneous nephrolithotomy, or extremely rare these days, open surgery, figure 4.156, an intravenous urogram, which will demonstrate the obstruction. Pinpoint the exact level of the stone is currently less often used because access to low-dose CT cup has increased. Figure 4.156 low-dose axial CT of urinary tract CT cup displays stone in left renal pelvis. In the clinic, urinary tract cancer. Most tumors that arise in the kidney are renal cell carcinomas. These tumors develop from the proximal tubular epithelium. Approximately 5% of tumors within the kidney are transitional cell tumors, which arise from the urothelium of the renal pelvis. Most patients typically have blood in the urine, hematuria, pain in the infrascapular region, loin, and a mass. Renal cell tumors, FIGS 4.157 and 4.158, are unusual because not only do they grow outward from the kidney, invading the fat and fascia, but they also spread into the renal vein. This venous extension is rare for any other type of tumor. So when seen, renal cell carcinoma should be suspected. In addition, the tumor may spread along the renal vein and into the inferior vena cava, and in rare cases can grow into the right atrium across the tricuspid valve and into the pulmonary artery. Treatment for most renal cancers is surgical removal, even when metastatic spread is present, because some patients show regression of metastases. Transitional cell carcinoma arises from the urothelium. The urothelium is present from the calyces to the urethra and behaves as a single unit. Therefore, when patients develop transitional carcinomas within the bladder, similar tumors, figure 4.157 tumor in the right kidney growing toward and possibly invading the duodenum, computed tomogram in the axial plane, may also be present within upper parts of the urinary tract. In patients with bladder cancer, the whole of the urinary tract must always be investigated to exclude the possibility of other tumors, figure 4.159. This is currently achieved by performing a dual-phase CT urogram that allows visualization of the renal parenchyma and the collecting system at the same time. Figure 4.158 tumor in the right kidney spreading into the right renal vein. Computed tomogram in the axial plane. Figure 4.159 transitional cell carcinoma in the pelvis of the right kidney. Coronal computed tomogram reconstruction. In the clinic, nephrostomy. A nephrostomy is a procedure where a tube is placed through the lateral or posterior abdominal wall into the renal cortex to lie within the renal pelvis. The function of this tube is to allow drainage of urine from the renal pelvis through the tube externally, figure 4.160. The kidneys are situated on the posterior abdominal wall, and in thin, healthy subjects may be only up to 2 to 3 centimeters from the skin. Access to the kidney is relatively straightforward because the kidney can be easily visualized under ultrasound guidance. Using local anesthetic, a needle can be placed under ultrasound direction through the skin into the renal cortex and into the renal pelvis. A series of wires and tubes can be passed through the needle to position the drainage catheter. The indications for such a procedure are many. In patients with distal ureteric obstruction, the back pressure of urine within the ureters and the kidney significantly impairs the function of the kidney. This will produce renal failure and ultimately death. Furthermore, a dilated obstructed system is also susceptible to infection. In many cases, there is not only obstruction producing renal failure, but also infected urine within the system. This radiograph demonstrates a double J stent antero-posterior view. The superior aspect of the double J stent is situated within the renal pelvis. The stent passes through the ureter. Describing the path of the ureter, and the tip of the double J stent is projected over the bladder, which appears as a slightly dense area on the radiograph. In the clinic, kidney transplant. Renal transplantation is now a common procedure undertaken in patients with end-stage renal failure. Transplant kidneys are obtained from either living or deceased donors. The living donors are carefully assessed because harvesting a kidney from a normal, healthy individual, even with modern-day medicine, carries a small risk. Deceased kidney donors are brain dead or have suffered cardiac death. The donor kidney is harvested with a small cuff of aortic and venous tissue. The ureter is also harvested. An ideal place to situate the transplant kidney is in the left or the right iliac fossa, figure 4.161. A curvilinear incision is made paralleling the iliac crest and pubic symphysis. The external oblique muscle, internal oblique muscle, transversus abdominis muscle, and transversalis fascia are divided. The surgeon identifies the parietal peritoneum but does not enter the peritoneal cavity. The parietal peritoneum is immediately retracted to reveal the external iliac artery, external. Abdominal aorta, common iliac artery. The left external iliac artery has been used to connect to the donor kidney, iliac vein, and bladder. In some instances, the internal iliac artery of the recipient is mobilized and anastomosed directly as an end-to-end procedure onto the renal artery of the donor kidney. Similarly, the internal iliac vein is anastomosed to the donor vein. In the presence of a small aortic cuff of tissue, the donor artery is anastomosed to the recipient external iliac artery, and similarly for the venous anastomosis. The ureter is easily tunneled obliquely through the bladder wall with a straightforward anastomosis. The left and right iliac fossae are ideal locations for the transplant kidney because a new space can be created without compromise to other structures. The great advantage of this procedure is the proximity to the anterior abdominal wall, which permits easy ultrasound visualization of the kidney and Doppler vascular assessment. Furthermore, in this position, biopsies are easily obtained. The extraperitoneal approach enables patients to make a swift recovery. Figure 4.161 kidney transplant A. This image demonstrates a Mr. angiogram of the bifurcation of the aorta. Attaching to the left external iliac artery is the donor artery for a kidney that has been transplanted into the left iliac fossa. B. Abdominal computed tomogram in the axial plane showing the transplanted kidney in the left iliac fossa. In the clinic, investigation of the urinary tract. After an appropriate history and examination of the patient, including a digital rectal examination to assess the prostate in men, special investigations are required. Cystoscopy. Cystoscopy is a technique that allows visualization of the urinary bladder and urethra using an optical system attached to a flexible or rigid tube. Cystoscope. Images are displayed on a monitor, as done in other endoscopic studies. Biopsies, bladder stone removal, removal of foreign bodies from the bladder, and bleeding cauterization can be performed during cystoscopy. Cystoscopy is helpful in establishing the causes of macroscopic and microscopic hematuria, assessing bladder and urethral diverticula and fistulas, as well as serving as a tool to investigate patients with voiding problems. EVU, intravenous urogram. An IVU is one of the most important and commonly carried out radiological investigations. Figure 4.162. The patient is injected with iodinated contrast medium. Most contrast media contain 3 iodine atoms spaced around a benzene ring. The relatively high atomic number of iodine compared to the atomic number of carbon, hydrogen, and oxygen attenuates the radiation beam. After intravenous injection, contrast media are excreted predominantly by glomerular filtration, although some are secreted by the renal tubules. This allows visualization of the collecting system as well as the ureters and bladder. Ultrasound. Ultrasound can be used to assess kidney size and the size of the calyces, which may be dilated when obstructed. Although the ureters are poorly visualized using ultrasound, the bladder can be easily seen when full. Ultrasound. Figure 4.162 coronal view of 3D urogram using multi-detector computed tomography. Measurements of bladder volume can be obtained before and after micturition. Nuclear medicine. Nuclear medicine is an extremely useful tool for investigating the urinary tract because radioisotope compounds can be used to estimate renal cell mass and function and assess the parenchyma for renal scarring. These tests are often very useful in children when renal scarring and reflux disease is suspected. Suprarenal glands. The suprarenal glands are associated with the superior pole of each kidney, figure 4.163. They consist of an outer cortex and an inner medulla. The right gland is shaped like a pyramid, whereas the left gland is semilunar in shape and the larger of the two. Anterior to the right suprarenal gland is part of the right lobe of the liver in the inferior vena cava, whereas anterior to the left suprarenal gland is part of the stomach, pancreas, and on occasion, the spleen. Parts of the diaphragm are posterior to both glands. The suprarenal glands are surrounded by the perinephric fat and enclosed in the renal fascia, though a thin septum separates each gland from its associated kidney. Suprarenal vasculature. The arterial supply to the suprarenal glands is extensive and arises from three primary sources, figure 4.163, as the bilateral inferior phrenic arteries pass upward from the abdominal aorta to the diaphragm. They give off multiple branches, superior suprarenal arteries to the suprarenal glands. A middle branch, middle suprarenal artery to the suprarenal glands usually arises directly from the abdominal aorta. Inferior branches, inferior suprarenal arteries from the renal arteries pass upward to the suprarenal glands. In contrast to this multiple arterial supply is the venous drainage, which usually consists of a single vein leaving the hilum of each gland. On the right side, the right suprarenal vein is short and almost immediately enters the inferior vena cava, while on the left side, the left suprarenal vein passes inferiorly to enter the left renal vein. Suprarenal innervation. The suprarenal gland is mainly innervated by preganglionic sympathetic fibers from spinal levels T8L1 that pass through both the sympathetic trunk and the prevertebral plexus without synapsing. These preganglionic fibers directly innervate cells of the adrenal medulla. Vasculature. Abdominal aorta. The abdominal aorta begins at the aortic hiatus of the diaphragm as a midline structure at approximately the lower level of vertebrates II, figure 4.164. It passes downward on the anterior surface of the bodies of vertebrae to live, ending just to the left of midline at the lower level of vertebra live. At this point, it divides into the right and left common iliac arteries. This bifurcation can be visualized on the anterior abdominal wall as a point approximately 2.5 centimeters below the umbilicus, or even with a line extending between the highest points of the iliac crest. Abdomen. As the abdominal aorta passes through the posterior abdominal region, the prevertebral plexus of nerves and ganglia covers its anterior surface. It is also related to numerous other structures. Anterior to the abdominal aorta as it descends are the pancreas and splenic vein, the left renal vein, and the inferior part of the duodenum, when several left lumbar veins cross it posteriorly as they pass to the inferior vena cava. Then on its right side are the cisterna chyli, thoracic duct, azygos vein, right crus of the diaphragm, and the inferior vena cava. On its left side is the left crus of the diaphragm. Branches of the abdominal aorta, table 4.3, can be classified as visceral branches supplying organs, and posterior branches supplying the diaphragm or body wall, or interminal branches. Visceral branches. The visceral branches are either unpaired or paired vessels. The three unpaired visceral branches that arise from the anterior surface of the abdominal aorta, figure 4.164, are the celiac trunk, which supplies the abdominal foregut, the superior mesenteric artery, which supplies the abdominal midgut, and table 4.3 branches of the abdominal aorta. Then the inferior mesenteric artery, which supplies the abdominal hindgut. The paired visceral branches of the abdominal aorta, figure 4.164, include the middle suprarenal arteries, small lateral branches of the abdominal aorta arising just above the renal arteries that are part of the multiple vascular supply to the suprarenal gland. The renal arteries, lateral branches of the abdominal aorta that arise just inferior to the origin of the superior mesenteric artery between vertebrae Lee and Lee, and supply the kidneys and the testicular or ovarian arteries, anterior branches of the abdominal aorta that arise below the origin of the renal arteries and pass downward and laterally on the anterior surface of the psoas major muscle. Posterior branches. The posterior branches of the abdominal aorta are vessels supplying the diaphragm or body wall. They consist of the inferior phrenic arteries, the lumbar arteries, and the median sacral artery, figure 4.164. Inferior phrenic arteries. The inferior phrenic arteries arise immediately inferior to the aortic hiatus of the diaphragm, either directly from the abdominal aorta as a common trunk from the abdominal aorta, or from the base of the celiac trunk, figure 4.164. Whatever their origin, they pass upward, provide some arterial supply to the suprarenal gland, and continue onto the inferior surface of the diaphragm. Artery branch origin part supplied celiac trunk anterior immediately inferior to the aortic hiatus of the abdominal. Foregut diaphragm superior mesenteric artery anterior immediately inferior to the celiac trunk abdominal. Midgut inferior mesenteric artery anterior, inferior to the renal arteries. Abdominal hindgut middle suprarenal arteries lateral, immediately superior to the renal arteries. Suprarenal glands renal arteries lateral, immediately inferior to the superior kidneys mesenteric artery testicular or ovarian arteries paired, anterior inferior to the renal arteries testes in male and ovaries in female. Inferior phrenic arteries lateral, immediately inferior to the aortic hiatus diaphragm lumbar arteries posterior, usually 4 pairs posterior abdominal wall, and spinal. Cord median sacral artery posterior, just superior to the aortic bifurcation, passes inferiorly across lumbar vertebrae, sacrum, and coccyx common iliac arteries. Terminal bifurcation usually occurs at the level of lip vertebra, lumbar arteries. There are usually 4 pairs of lumbar arteries arising from the posterior surface of the abdominal aorta, figure 4.64. They run laterally and posteriorly over the bodies of the lumbar vertebrae, continue laterally, passing posterior to the sympathetic trunks and between the transverse processes of adjacent lumbar vertebrae, and reach the abdominal wall. From this point onward, they demonstrate a branching pattern similar to a posterior intercostal. In the clinic, abdominal aortic stent graft. An abdominal aortic aneurysm is a dilation of the aorta, and generally tends to occur in the infrarenal region, the region at or below the renal arteries. As the aorta expands, the risk of rupture increases, and it is now generally accepted that when an aneurysm reaches 5.5 centimeters or greater, an operation will significantly benefit the patient. With the aging population, the number of abdominal aortic aneurysms is increasing. Moreover, with the increasing use of imaging techniques, a number of abdominal aortic aneurysms are identified in asymptomatic patients. For many years, the standard treatment for repair was an open operative technique, which involved a large incision from the xiphoid process of the sternum to the symphysis pubis and dissection of the aneurysm. The aneurysm was excised and a tubular woven graft was sewn into place. Recovery may take a number of days, even weeks, and most patients would be placed in the intensive care unit after the operation. artery, which includes providing segmental branches that supply the spinal cord. Median sacral artery. The final posterior branch is the median sacral artery, figure 4.164. This vessel arises from the posterior surface of the abdominal aorta, just superior to the bifurcation, and passes in an inferior direction. First over the anterior surface of the lower lumbar vertebrae, and then over the anterior surface of the sacrum and coccyx. Further developments and techniques have led to a new type of procedure being performed to treat abdominal aortic aneurysms, the endovascular graft, figure 4.165. The technique involves surgically dissecting the femoral artery below the inguinal ligament. A small incision is made in the femoral artery, and the preloaded compressed graft with metal support struts is passed on a large catheter into the abdominal aorta through the femoral artery. Using X-ray for guidance, the graft is opened, lining the inside of the aorta. Limb attachments are made to the graft that extend into the common iliac vessels. This bifurcated tube device effectively excludes the abdominal aortic aneurysm. This type of device is not suitable for all patients. Patients who receive this device do not need to go to the intensive care unit. Many patients leave the hospital within 24 to 48 hours. Importantly, this device can be used for patients who are deemed unfit for open surgical repair. Figure 4.165, volume rendered reconstruction using multi-detector computed tomography of patient with an infrarenal abdominal aortic aneurysm before A and after B endovascular aneurysm repair. Note the image only demonstrates the intraluminal contrast and not the entire vessel. White patches in the aorta represent intramural calcium, inferior vena cava. The inferior vena cava returns blood from all structures below the diaphragm to the right atrium of the heart. It is formed when the two common iliac veins come together at the level of vertebra LV, just to the right of midline. It ascends through the posterior abdominal region anterior to the vertebral column immediately to the right of the abdominal aorta. Figure 4.166 continues in a superior direction and leaves the abdomen by piercing the central tendon of the diaphragm at the level of vertebra TVI. During its course, the anterior surface of the inferior vena cava is crossed by the right common iliac artery, the root of the mesentery, the right testicular or ovarian artery, the inferior part of the duodenum, the head of the pancreas, the superior part, the duodenum, the bile duct, the portal vein, and the liver, which overlaps and on occasion completely surrounds the vena cava. Figure 4.66. Tributaries to the inferior vena cava include the common iliac veins, the lumbar veins, right testicular or ovarian vein, and renal veins, right suprarenal vein, inferior phrenic veins, and hepatic veins. There are no tributaries from the abdominal part of the gastrointestinal tract, the spleen, the pancreas, or the gallbladder, because veins from these structures are components of the portal venous system, which first passes through the liver. Of the venous tributaries mentioned above, the lumbar veins are unique in their connections and deserve special attention. Not all of the lumbar veins drain directly into the inferior vena cava. Figure 4.167. The fifth lumbar vein generally drains into the iliolumbar vein, a tributary of the common iliac vein. The third and fourth lumbar veins usually drain into the inferior vena cava. The first and second lumbar veins may empty into the ascending lumbar veins. The ascending lumbar veins are long anastomosing venous channels that connect the common iliac, iliolumbar, and lumbar veins with the azygos and hemiazygos veins of the thorax. Figure 4.167. If the inferior vena cava becomes blocked, the ascending lumbar veins become important collateral channels between the lower and upper parts of the body. In the clinic, inferior vena cava filter. Deep vein thrombosis is a potentially fatal condition where a clot thrombus is formed in the deep venous system of the legs and the veins of the pelvis. Virchow described the reasons for thrombus formation as decreased blood flow, abnormality of the constituents of blood, and abnormalities of the vessel wall. Common predisposing factors include hospitalization and surgery, the oral contraceptive pill, smoking, and air travel. Other factors include clotting abnormalities, e.g., protein S and protein C deficiency. The diagnosis of deep vein thrombosis may be difficult to establish, with symptoms including leg swelling and pain and discomfort in the calf. It may also be an incidental finding. In practice, patients with suspected deep vein thrombosis undergo a D-dimer blood test, which measures levels of a fibrin degradation product. If this is positive, there is a high association with deep vein thrombosis. The consequences of deep vein thrombosis are twofold. Occasionally, the clot may dislodge and pass into the venous system through the right side of the heart and into the main pulmonary arteries. If the clots are of significant size, they obstruct blood flow to the lung and may produce instantaneous death. Secondary complications include destruction of the normal valvular system in the legs, which may lead to venous incompetency and chronic leg swelling with ulceration. The treatment for deep vein thrombosis is prevention. In order to prevent deep vein thrombosis, patients are optimized by removing all potential risk factors. Subcutaneous heparin may be injected, and the patient wears compression stockings to prevent venous stasis while in the hospital. In certain situations, it is not possible to optimize the patient with prophylactic treatment, and it may be necessary to insert a filter into the inferior vena cava that traps any large clots. It may be removed after the risk period has ended. Lymphatic system. Lymphatic drainage for most deep structures and regions of the body below the diaphragm converges mainly on collections of lymph nodes and vessels associated with the major blood vessels of the posterior abdominal region, figure 4.168. The lymph then predominantly drains into the thoracic duct. Major lymphatic channels that drain different regions of the body as a whole are summarized in Table 4.4. Also see Chapter 1 pp. 27 to 28 for discussion of lymphatics in general. Pre-aortic and lateral aortic or lumbar nodes, para-aortic nodes, approaching the aortic bifurcation. The collections of lymphatics associated with the two common iliac arteries and veins merge, and multiple groups of lymphatic vessels and nodes associated with the abdominal aorta and inferior. Figure 4.168 Abdominal lymphatics. Table 4.4 Lymphatic drainage. Vena cava pass superiorly. These collections may be subdivided into pre-aortic nodes, which are anterior to the abdominal aorta, and right and left lateral aortic or lumbar nodes, para-aortic nodes, which are positioned on either side of the abdominal aorta. Figure 4.168. As these collections of lymphatics pass through the posterior abdominal region, they continue to collect lymph from a variety of structures. The lateral aortic or lumbar lymph nodes, para-aortic nodes, receive lymphatics from the body wall, the kidneys, the suprarenal glands, and the testes or ovaries. The pre-aortic nodes are organized around the three interior branches of the abdominal aorta that supply the in-the-clinic retroperitoneal lymph node surgery. From a clinical perspective, retroperitoneal lymph nodes are arranged in two groups. The pre-aortic lymph node group drains lymph from the embryological midline structures such as the liver, bowel, and pancreas. The para-aortic lymph node group, the lateral aortic or lumbar nodes, on either side of the aorta, drain lymph from bilateral structures such as the kidneys and adrenal glands. Organs embryologically derived from the posterior abdominal wall also drain lymph to these nodes. These organs include the ovaries and the testes. Importantly, the testes do not drain lymph to the inguinal regions. In general, lymphatic drainage follows standard predictable routes. However, in the presence of disease, alternate routes of lymphatic drainage will occur. There are a number of causes for enlarged retroperitoneal lymph nodes. In the adult, massively enlarged lymph nodes are a feature of lymphoma, and smaller lymph node enlargement is observed in the presence of infection and metastatic malignant spread of disease, e.g., colon cancer. The treatment for malignant lymph node disease is based upon a number of factors, including the site of the primary tumor, e.g., bowel, and its histological cell type. Normally, the primary tumor is surgically removed and the lymph node spread and metastatic organ spread, e.g., to the liver and the lungs, are often treated with chemotherapy and radiotherapy. Abdominal part of the gastrointestinal tract, as well as the spleen, pancreas, gallbladder, and liver, they are divided into celiac, superior mesenteric, and inferior mesenteric nodes and receive lymph from the organ supplied by the similarly named arteries. Finally, the lateral aortic or lumbar nodes form the right and left lumbar trunks, whereas the pre-aortic nodes form the intestinal trunk, figure 4.168. These trunks come together and form a confluence that at times appears as a saccular dilation, the cisterna chyli. This confluence of lymph trunks is posterior to the right side of the abdominal aorta and anterior to the bodies of vertebrae Lee and Lehigh. It marks the beginning of the thoracic duct. In certain instances, it may be considered appropriate to resect the lymph nodes in the retroperitoneum, e.g., for testicular cancer. The surgical approach to retroperitoneal lymph node resection involves a lateral paramedian incision in the midclavicular line. The three layers of the anterolateral abdominal wall, external oblique, internal oblique, and transversus abdominis are opened, and the transversalis fascia is divided. The next structure the surgeon sees is the parietal peritoneum. Instead of entering the parietal peritoneum, which is standard procedure for most intra-abdominal operations, the surgeon gently pushes the parietal peritoneum toward the midline, which moves the intra-abdominal contents and allows a clear view of the retroperitoneal structures. On the left, the para-aortic lymph node group is easily demonstrated, with a clear view of the abdominal aorta and kidney. On the right, the inferior vena cava is demonstrated and has to be retracted to access the right para-aortic lymph node. The next structure the surgeon sees is the parietal peritoneum. Instead of entering the parietal peritoneum, which is standard procedure for most intra-abdominal operations, the surgeon gently pushes the parietal peritoneum toward the midline, which moves the intra-abdominal contents and allows a clear view of the retroperitoneal structures. On the left, the para-aortic lymph node group is easily demonstrated, with a clear view of the abdominal aorta and kidney. On the right, the inferior vena cava is demonstrated and has to be retracted to access the right para-aortic lymph node chain. The procedure of retroperitoneal lymph node dissection is extremely well tolerated and lacks the problems of entering the peritoneal cavity, e.g. paralytic ileus. Unfortunately, a complication of a vertical incision in the midclavicular line is division of the segmental nerve supply to the rectus abdominis muscle. This produces muscle atrophy and asymmetrical proportions of the anterior abdominal wall, nervous system in the posterior abdominal region. Several important components of the nervous system are in the posterior abdominal region. These include the sympathetic trunks and associated splanchnic nerves, the plexus of nerves and ganglia associated with the abdominal aorta, and the lumbar plexus of nerves, sympathetic trunks and splanchnic nerves. The sympathetic trunks pass through the posterior abdominal region anterolateral to the lumbar vertebral bodies before continuing across the sacral promontory and into the pelvic cavity, figure 4.169. Along their course, small raised areas are visible. These represent collections of neuronal cell bodies, primarily postganglionic neuronal cell bodies, which are located outside the central nervous system. They are sympathetic paravertebral ganglia. There are usually 4 ganglia along the sympathetic trunks in the posterior abdominal region. Also associated with the sympathetic trunks in the posterior abdominal region are the lumbar splanchnic nerves, figure 4.169. These components of the nervous system pass from the sympathetic trunks to the plexus of nerves and ganglia associated with the abdominal aorta. Usually 2 to 4 lumbar splanchnic nerves carry preganglionic sympathetic fibers and visceral afferent fibers. Figure 4.169 sympathetic trunks passing through the posterior abdominal region. Abdominal prevertebral plexus and ganglia. The abdominal prevertebral plexus is a network of nerve fibers surrounding the abdominal aorta. It extends from the aortic hiatus of the diaphragm to the bifurcation of the aorta into the right and left common iliac arteries. Along its route, it is subdivided into smaller, named plexuses Fig 4170, beginning at the diaphragm and moving inferiorly. The initial accumulation of nerve fibers is referred to as the celiac plexus. This subdivision includes nerve fibers associated with the roots of the celiac trunk and superior mesenteric artery. Continuing inferiorly, the plexus of nerve fibers extending from just below the superior mesenteric artery to the aortic bifurcation is the abdominal aortic plexus, figure 4.170. At the bifurcation of the abdominal aorta, the abdominal prevertebral plexus continues inferiorly as the superior hypogastric plexus. Throughout its length, the abdominal prevertebral plexus is a conduit for in preganglionic sympathetic and visceral afferent fibers from the thoracic and lumbar splanchnic nerves, preganglionic parasympathetic and visceral afferent fibers from the vagus nerves X, and triganglionic parasympathetic fibers from the pelvic splanchnic nerves, figure 4.171. Associated with the abdominal prevertebral plexus are clumps of nervous tissue, the prevertebral ganglia, which are collections of postganglionic sympathetic neuronal cell bodies in recognizable aggregations along the abdominal prevertebral plexus. They are usually named after the nearest branch of the abdominal aorta. They are therefore referred to as celiac. Superior mesenteric aortocarinal and inferior mesenteric ganglia, figure 4.172. These structures, along with the abdominal prevertebral plexus, play a critical role in the innervation of the abdominal viscera. Common sites for pain referred from the abdominal viscera and from the heart are given in Table 4.5, figure 4.172, prevertebral ganglia associated with the prevertebral plexus. Table 4.5, referred pain pathways, visceral afferents, organ heart foregut, organs supplied by celiac trunk, midgut organs supplied by superior mesenteric artery, kidneys, and upper ureter hindgut, organs supplied by inferior mesenteric artery and lower ureter afferent pathway, thoracic splanchnic nerves, greater splanchnic nerve, lesser splanchnic nerve, least splanchnic nerve, lumbar splanchnic nerve, spinal cord, level T1 to T4, T5 to T9, or T10, T9, T10, or T10, T11, T12, L1, L2, referral area, upper thorax and medial arm, lower thorax and epigastric region, umbilical region, flanks, lateral regions, pubic region, lateral and anterior thighs and groin, lumbar plexus. The lumbar plexus is formed by the anterior rami of nerves L1 to L3 and most of the anterior ramus of L4, figure 4.173 and table 4.6. It also receives a contribution from the T12 subcostal nerve. Branches of the lumbar plexus include the iliohypogastric, ilioinguinal, and genitofemoral nerves, the lateral cutaneous nerve of the thigh, lateral femoral cutaneous, and femoral and obturator nerves. The lumbar plexus forms in the substance of the psoas major muscle anterior to its attachment to the transverse processes of the lumbar vertebrae, Fig 4. Therefore, relative to the psoas major muscle, the various branches emerge either anterior genitofemoral nerve, and medial obturator nerve, or lateral iliohypogastric, ilioinguinal, and femoral nerves, and the lateral cutaneous nerve of the thigh, iliohypogastric and ilioinguinal nerves L1. The iliohypogastric and ilioinguinal nerves arise as a single trunk from the anterior ramus of nerve L1, figure 4.1, either before or soon after emerging from the lateral border of the psoas major muscle. This single trunk divides into the iliohypogastric and the ilioinguinal nerves. Table 4.6 branches of the lumbar plexus branch, iliohypogastric, ilioinguinal, genitofemoral, lateral cutaneous nerve of thigh obturator, femoral origin, anterior ramus L1, anterior ramus L1, anterior rami L1 and L2, anterior rami L2 and L3, anterior rami L2 to L4, anterior rami L2 to L4, spinal segments L1, 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 L2, L2, L3, L2 to L4, L2 to L4 function. Motor internal oblique and transversus abdominis internal oblique and transversus abdominis genital branch. Male cremasteric muscle obturator externus, pectinus, and muscles in medial compartment of thigh iliacus, pectinus, and muscles in anterior compartment of thigh function. Sensory posterolateral gluteal skin and skin in pubic region, skin in the upper medial thigh, and either the skin over the root of the penis and anterior scrotum or the mons. Pubis and labium majus genital branch, skin of anterior scrotum or skin of mons pubis and labium majus femoral branch, skin of upper anterior, thigh skin on anterior and lateral thigh to the knee skin on medial aspect of the thigh skin on anterior thigh and medial surface of leg, iliohypogastric nerve. The iliohypogastric nerve passes across the anterior surface of the quadratus lumborum muscle, posterior to the kidney. It pierces the transversus abdominis muscle and continues anteriorly around the body between the transversus abdominis and internal oblique muscles. Above the iliac crest, a lateral cutaneous branch pierces the internal and external oblique muscles to supply the posterolateral gluteal skin, figure 4.175. The remaining part of the iliohypogastric nerve, the anterior cutaneous branch, continues in an anterior direction, piercing the internal oblique, just medial to the anterior superior iliac spine, as it continues in an obliquely downward and medial direction, becoming cutaneous just above the superficial inguinal ring. After piercing the aponeurosis of the external oblique, it distributes to the skin in the pubic region, figure 4.175. Throughout its course, it also supplies branches to the abdominal musculature. Ilioinguinal nerve. The ilioinguinal nerve is smaller than and inferior to the iliohypogastric nerve as it crosses the quadratus lumborum muscle. Its course is more oblique than that of the iliohypogastric nerve, and it usually crosses part of the iliacus muscle on its way to the iliac crest. Near the anterior end of the iliac crest, it pierces the transversus abdominis muscle, and then pierces the internal oblique muscle and enters the inguinal canal. The ilioinguinal nerve emerges through the superficial inguinal ring along with the spermatic cord and provides cutaneous innervation to the upper medial thigh, the root of the penis, and the anterior surface of the scrotum in men, or the mons pubis and labia majus in women, fig 4.175. Throughout its course, it also supplies branches to the abdominal musculature, genitofemoral nerve L1 and L2. The genitofemoral nerve arises from the anterior rami of nerves L1 and L2, figure 4.173. It passes downward in the substance of the psoas major muscle until it emerges on the anterior surface of the psoas major. It then descends on the surface of the muscle in a retroperitoneal position, passing posterior to the ureter. It eventually divides into genital and femoral branches. The genital branch continues downward and enters the inguinal canal through the deep inguinal ring. It continues through the canal and, in men, innervates the cremasteric muscle and terminates on the skin in the upper anterior part of the scrotum and In women, accompanies the round ligament of the uterus and terminates on the skin of the mons pubis and labia majus. The femoral branch descends on the lateral side of the external iliac artery and passes posterior to the inguinal ligament, entering the femoral sheath lateral to the femoral artery. It pierces the anterior layer of the femoral sheath and the fascia lata to supply the skin of the upper anterior thigh, Fig. 4175, lateral cutaneous nerve of thigh L2 and L3. The lateral cutaneous nerve of the thigh arises from the anterior rami of nerves L2 and L3, Fig. 473. It emerges from the lateral border of the psoas major muscle, passing obliquely downward across the iliacus muscle toward the anterior superior iliac spine, Fig. 475. It passes posterior to the inguinal ligament and enters the thigh. The lateral cutaneous nerve of the thigh supplies the skin on the anterior and lateral thigh to the level of the knee, Fig. 4175. Obturator nerve L2 to L4. The obturator nerve arises from the anterior rami of nerves L2 to L4, Figure 4117. It descends in the psoas major muscle, emerging from its medial side near the pelvic brim, Figure 4.174. The obturator nerve continues posterior to the common iliac vessels, passes across the lateral wall of the pelvic cavity, and enters the obturator canal, through which the obturator nerve gains access to the medial compartment of the thigh. In the area of the obturator canal, the obturator nerve divides into anterior and posterior branches. On entering the medial compartment of the thigh, the two branches are separated by the obturator externus and adductor brevis muscles. Throughout their course through the medial compartment, these two branches supply articular branches to the hip joint and muscular branches to the obturator externus, pectinis, adductor longus, gracilis, adductor brevis, and adductor magnus muscles. In association, cutaneous branches to the medial aspect of the thigh, and, in association with the saphenous nerve, cutaneous branches to the medial aspect of the upper part of the leg, and articular branches to the knee joint, Fig, and articular branches femoral nerve L2 to L4. The femoral nerve arises from the anterior rami of nerves L2 to L4, Fig. 4.173. It descends through the substance of the psoas major muscle, emerging from the lower lateral border of the psoas major, Fig. 4.174. Continuing its descent, the femoral nerve lies between the lateral border of the psoas major and the anterior surface of the iliacus muscle. It is deep to the iliacus fascia and lateral to the femoral artery as it passes posterior to the inguinal ligament and enters the anterior compartment of the thigh. Upon entering the thigh, it immediately divides into multiple branches. Cutaneous branches of the femoral nerve include a medial and intermediate cutaneous nerves supplying the skin on the anterior surface of the thigh, and the saphenous nerve supplying the skin on the medial surface of the leg, Figure 4.175. Muscular branches innervate the iliacus, pectinus, sartorius, rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis muscles. Articular branches supply the hip and knee joints. Surface anatomy. Abdomen surface anatomy. Visualization of the position of abdominal viscera is fundamental to a physical examination. Some of these viscera, or their parts, can be felt by palpating through the abdominal wall. Surface features can be used to establish the positions of deep structures, defining the surface projection of the abdomen. Palpable landmarks can be used to delineate the extent of the abdomen on the surface of the body. These landmarks are the costal margin above and the pubic tubercle, anterior superior iliac spine, and iliac crest below, Figure 4.176. The costal margin is readily palpable and separates the abdominal wall from the thoracic wall. A line between the anterior superior iliac spine and the pubic tubercle marks the position of the inguinal ligament, which separates the anterior abdominal wall above from the thigh of the lower limb below. The iliac crest separates the posterolateral abdominal wall from the gluteal region of the lower limb. The upper part of the abdominal cavity projects above the costal margin to the diaphragm, and therefore abdominal viscera in this region of the abdomen are protected by the thoracic wall. The level of the diaphragm varies during the breathing cycle. The dome of the diaphragm on the right can reach as high as the fourth costal cartilage during forced expiration. Diaphragm are indicated. How to find the superficial inguinal ring. The superficial inguinal ring is an elongate triangular defect in the aponeurosis of the external oblique, Fig. 4.177. It lies in the lower medial aspect of the anterior abdominal wall and is the external opening of the inguinal canal. The inguinal canal and superficial ring are larger in men than in women. In men, structures that pass between the abdomen and the testis pass through the inguinal canal and superficial inguinal ring. Figure 4.177 groin, A in a man, B in a woman. C. Examination of the superficial inguinal ring and related regions of the inguinal canal in a man. Abdomen. In women, the round ligament of the uterus passes through the inguinal canal and superficial inguinal ring to merge with connective tissue above the labium majus. The superficial inguinal ring is superior to the pubic crest and tubercle and to the medial end of the inguinal ligament. In men, the superficial inguinal ring can be easily located by following the spermatic cord superiorly to the lower abdominal wall. The external spermatic fascia of the spermatic cord is continuous with the margins of the superficial inguinal ring. In women, the pubic tubercle can be palpated and the ring is superior and lateral to it. The deep inguinal ring, which is the internal opening to the inguinal canal, lies superior to the inguinal ligament, midway between the anterior superior iliac spine and pubic symphysis. The pulse of the femoral artery can be felt in the same position but below the inguinal ligament, because the superficial inguinal ring is the site where inguinal hernias appear, particularly in men. The ring and related parts of the inguinal canal are often evaluated during physical examination. How to determine lumbar vertebral levels. Lumbar vertebral levels are useful for visualizing the positions of viscera and major blood vessels. The approximate positions of the lumbar vertebrae can be established using palpable or visible landmarks. Fig. 41178. A horizontal plane passes through the medial ends of the ninth costal cartilages in the body of the live vertebra. This transpyloric plane cuts through the body midway between the suprasternal jugular notch and the pubic symphysis. Fig. 4.178. Landmarks used for establishing the positions of lumbar vertebrae are indicated. Anterior view of the abdominal region of a man. A horizontal plane passes through the lower edge of the costal margin, 10th costal cartilage, and the body of the levae vertebra. The umbilicus is normally on a horizontal plane that passes through the disc between the levae and levae vertebrae. A horizontal plane, supracristal plane, through the highest point on the iliac crest passes through the spine and body of the levae vertebra. A plane through the tubercles of the crest of the ilium passes through the body of the LV vertebra. Visualizing structures at the LI vertebral level. The LI vertebral level is marked by the transpyloric plane, which cuts transversely through the body midway between the jugular notch and pubic symphysis and through the ends of the ninth costal cartilages. Figure 4.179. At this level are the beginning and upper limit of the end of the duodenum, the ela of the kidneys, the neck of the back of the pancreas, and the origin of the superior mesenteric artery from the aorta. The left and right colic flexures also are close to this level. Fig. 4.179I vertebral level, and the important viscera associated with this level. Anterior view of the abdominal region of a man, visualizing the position of major blood vessels. Each of the vertebral levels in the abdomen is related to the origin of major blood vessels. Figure 4.180. The celiac trunk originates from the aorta at the upper border of the levae vertebra, when the superior mesenteric artery originates at the lower border of the levae vertebra. The renal arteries originate at approximately the lee vertebra. The inferior mesenteric artery originates at the lee vertebra. The aorta bifurcates into the right and left common iliac arteries at the level of the left vertebra. Left and right common iliac veins join to form the inferior vena cava at the LV vertebral level, using abdominal quadrants to locate major viscera. The abdomen can be divided into quadrants by a vertical median plane and a horizontal transumbilical plane, which passes through the umbilicus, figure 4.181, and the liver and gallbladder are in the right upper quadrant, and the stomach and spleen are in the left upper quadrant. The cecum and appendix are in the right lower quadrant. The end of the descending colon and sigmoid colon are in the left lower quadrant. Most of the liver is under the right dome of the diaphragm and is deep to the lower thoracic wall. The inferior margin of the liver can be palpated descending below the right costal margin when a patient is asked to inhale deeply. On deep inspiration, the edge of the liver can be felt slipping under the palpating fingers placed under the costal margin. A common surface projection of the appendix is McBurney's point, which is 1/3 of the way up along a line from the right anterior superior iliac spine to the umbilicus. Fig. 4.181. Abdominal quadrants and the positions of major viscera, interior view of a man, defining surface regions to which pain from the gut is referred. The abdomen can be divided into 9 regions by a midclavicular sagittal plane on each side, and by the subcostal and intertubercular planes, which pass through the body transversely, fig. 40 transversely. These planes separate the abdomen into 3 central regions: epigastric, umbilical, pubic, and regions on each side: hypochondrium, flank, groin. Pain from the abdominal part of the foregut is referred to the epigastric region. Pain from the midgut is referred to the umbilical region, and pain from the hindgut is referred to the pubic region. Where to find the kidneys? The kidneys project onto the back on either side of the midline and are related to the lower ribs, figure 4.183. And the left kidney is a little higher than the right and reaches as high as rib G, and the superior pole of the right kidney reaches only as high as rib swell. The lower poles of the kidneys occur around the level of the disc between the lie and lip vertebrae. The ela of the kidneys and the beginnings of the ureters are at approximately the lay vertebra. The ureters descend vertically anterior to the tips of the transverse processes of the lower lumbar vertebrae and enter the pelvis. Where to find the spleen? The spleen projects onto the left side and back in the area of ribs 9 to she, figure 4.184. The spleen follows the contour of rib X and extends from the superior pole of the left kidney to just posterior to the mid-axillary line. Figure 4.183, surface projection of the kidneys and ureters. Posterior view of the abdominal region of a woman. Figure 4.184, surface projection of the spleen. Posterior view of a man. Clinical cases. Case 1. Traumatic rupture of the diaphragm. A 45-year-old man had mild epigastric pain, and a diagnosis of esophageal reflux was made. He was given appropriate medication, which worked well. However, at the time of the initial consultation, the family practitioner requested a chest radiograph, which demonstrated a prominent hump on the left side of the diaphragm and old rib fractures. The patient was recalled for further questioning. He was extremely pleased with the treatment he had been given for his gastroesophageal reflux, but was concerned about being recalled for further history and examination. During the interview, he revealed that he had previously been involved in a motorcycle accident and had undergone a laparotomy for a rupture. The patient did not recall what operation was performed, but was assured at the time that the operation was a great success. The patient is likely to have undergone a splenectomy. In any patient who has had severe blunt abdominal trauma, such as that caused by a motorcycle accident, lower left-sided rib fractures are an extremely important sign of appreciable trauma. A review of the patient's old notes revealed that at the time of the injury, the spleen was removed surgically, but it was not appreciated that there was a small rupture of the dome of the left hemidiaphragm. The patient gradually developed a hernia through which bowel could enter, producing the hump on the diaphragm seen on the chest radiograph. Because this injury occurred many years ago and the patient has been asymptomatic, it is unlikely that the patient will come to any harm and was discharged. Case 2. Chronic thrombosis of the inferior vena cava. A medical student was asked to inspect the abdomen of 2 patients. On the first patient, he noted irregular veins radiating from the umbilicus. On the second patient, he noted irregular veins coursing in a caudal to cranial direction over the anterior abdominal wall from the groin to the chest. He was asked to explain his findings and determine the significance of these features. In the first patient, the veins were draining radially away from the periumbilical region. In normal individuals, enlarged veins do not radiate from the umbilicus. In patients with portal hypertension, the portal venous pressure is increased as a result of hepatic disease. Small collateral veins develop at and around the obliterated umbilical vein. These veins pass through the umbilicus and drain onto the anterior abdominal wall, forming a portosystemic anastomosis. The eventual diagnosis for this patient was cirrhosis of the liver. The finding of veins draining in a caudal cranial direction on the anterior abdominal wall in the second patient is not typical for veins on the anterior abdominal wall. When veins are so prominent, it usually implies that there is an obstruction to the normal route of venous drainage and an alternative route has been taken. Typically, blood from the lower limbs and the retroperitoneal organs drains into the inferior vena cava and from here to the right atrium of the heart. This patient had a chronic thrombosis of the inferior vena cava, preventing blood from returning to the heart by the usual route. Blood from the lower limbs and the pelvis may drain via a series of collateral vessels, some of which include the superficial inferior epigastric veins, which run in the superficial fascia. These anastomose with the superior, superficial, and deep epigastric venous systems to drain into the internal thoracic veins, which in turn drain into the brachiocephalic veins and the superior vena cava. After the initial inferior vena cava thrombosis, the veins of the anterior abdominal wall and other collateral pathways hypertrophy to accommodate the increase in blood flow. Case 3. Carcinoma of the head of the pancreas. A 52-year-old woman visited her family physician with complaints of increasing lethargy and vomiting. The physician examined her and noted that, compared to previous visits, she had lost significant weight. She was also jaundiced, and on examination of the abdomen, a well-defined 10 cm rounded mass was palpable below the liver edge in the right upper quadrant. Figure 4 point up. The clinical diagnosis was carcinoma of the head of the pancreas. It is difficult to appreciate how such a precise diagnosis can be made clinically when only 3 clinical signs have been described. The patient's obstruction was in the distal bile duct. Figure 4.185 tumor in the head of the pancreas. Computed tomogram in the axial plane. When a patient has jaundice, the causes are excessive breakdown of red blood cells prehepatic, hepatic failure, hepatic jaundice, and posthepatic causes, which include obstruction along the length of the biliary tree. The patient had a mass in her right upper quadrant that was palpable below the liver. This was the gallbladder. In healthy individuals, the gallbladder is not palpable. An expanded gallbladder indicates obstruction either within the cystic duct or below the level of the cystic duct insertion, i.e. the bile duct. The patient's vomiting was related to the position of the tumor. It is not uncommon for vomiting and weight loss, cachexia, to occur in patients with a malignant disease. The head of the pancreas lies within the curve of the duodenum, primarily adjacent to the descending part of the duodenum. Any tumor mass in the region of the head of the pancreas is likely to expand and may encase and invade the duodenum. Unfortunately, in this patient's case, this happened, producing almost complete obstruction. Further discussion with the patient revealed that she was vomiting relatively undigested food soon after each meal. A CT scan demonstrated further complications. In the region of the head and neck of the pancreas are complex anatomical structures, which may be involved with a malignant process. The CT scan confirmed a mass, in the region of the head of the pancreas, which invaded the descending part of the duodenum. The mass extended into the neck of the pancreas and had blocked the distal part of the bile duct and the pancreatic duct. Posteriorly, the mass had directly invaded the portal venous confluence of the splenic and superior mesenteric veins, producing a series of gastric, splenic, and small bowel varices. This patient underwent palliative chemotherapy but died 7 months later. Case 4. Metastatic lesions in the liver. A 44-year-old woman had been recently diagnosed with melanoma on the toe and underwent a series of investigations. Melanoma, properly called malignant melanoma, can be an aggressive form of skin cancer that spreads to lymph nodes and multiple other organs throughout the body. The malignant potential is dependent upon its cellular configuration and also the depth of its penetration through the skin. The patient developed malignant melanoma in the foot, which spread to the lymph nodes of the groin. The inguinal lymph nodes were resected. However, it was noted on follow-up imaging that the patient had developed 2 metastatic lesions within the right lobe of the liver. Surgeons and physicians considered the possibility of removing these lesions. A CT scan was performed that demonstrated the lesions within segments V and VI of the liver Fig 4.186. The segmental anatomy of the liver is important because it enables the surgical planning for resection. The surgery was undertaken and involved identifying the portal vein and the confluence of the right and left hepatic ducts. The liver was divided in the imaginary principal plane of the middle hepatic vein. The main hepatic duct and biliary radicals were ligated, and the right liver was successfully resected. The segments remaining included the left lobe of the liver. The patient underwent a surgical resection of segments V5, 7, and V8. The remaining segments included IVA, IVB, I2, and 3. It is important to remember that the lobes of the liver do not correlate with the hepatic volume. The left lobe of the liver contains only segments 2 and 3. The right lobe of the liver contains segments I4, V, Vi, 7, and V8. Hence, cross-sectional imaging is important when planning surgical segmental resection. Fig 4.186. This post-contrast computed tomogram in the axial plane demonstrates 2 metastases situated within the right lobe of the liver. The left lobe of the liver is clear. The larger of the 2 metastases is situated to the right of the middle hepatic vein, which lies in the principal plane of the liver dividing the left and right sides of the liver. Case 5. Liver biopsy in patients with suspected liver cirrhosis. A 55-year-old man developed severe jaundice and a massively distended abdomen. A diagnosis of cirrhosis of the liver was made, and further confirmatory tests demonstrated that the patient had significant ascites, free fluid within the peritoneal cavity. A liver biopsy was necessary to confirm the cirrhosis, but there was some debate about how this biopsy should be obtained. EFIG 41187. In patients with cirrhosis, it is important to determine the extent of the cirrhosis and the etiology. History, examination, and blood tests are useful and are supported by complex radiological investigations. To begin treatment and determine the prognosis, a sample of liver tissue must be obtained. However, there are important issues to consider when taking a liver biopsy from a patient with suspected cirrhosis. One issue is liver function. EFIG 4.187 transjugular liver biopsy needle in the right hepatic vein. Radiograph. The liver function of patients with suspected liver disease is poor, as demonstrated by the patient's jaundice and inability to conjugate bilirubin. Importantly, because some liver products are blood clotting factors involved in the clotting cascade, the blood clotting ability of patients with severe liver disease is significantly impaired. These patients, therefore, have a high risk of bleeding. Another issue is the presence of ascites. Normally, the liver rests against the lateral and anterior abdominal walls. This direct contact can be useful for care after a liver biopsy has been obtained. After the procedure, the patient lies over the region where the biopsy has been obtained and the weight of the liver stems any localized bleeding. When patients have significant ascites, the liver cannot be compressed against the walls of the abdomen and blood may pour freely into the acidic fluid. The patient has ascites, so another approach for a liver biopsy must be considered. The patient was referred to the radiology department for a transjugular liver biopsy. The skin around the jugular vein in the neck was anesthetized. Access was obtained through insertion of a needle and a guide wire. The guide wire was advanced through the right internal jugular vein and into the right brachiocephalic vein. It entered the superior vena cava, was passed along the posterior wall of the atrium, and entered the superior aspect of the inferior vena cava. A catheter was inserted over the wire and directed into the right hepatic vein. Using a series of dilators, the hole was enlarged, and a biopsy needle was placed over the wire and into the right hepatic vein. The liver was biopsied through the right hepatic vein, and the biopsy sample was removed. A simple suture was used to close the internal jugular vein in the neck, and minor compression stemmed any blood flow. Assuming that the biopsy needle does not penetrate the liver capsule, it is not important how much the patient bleeds from the liver, because this bleeding will enter the hepatic vein and is immediately returned to the circulation. Case 6. Hodgkin's lymphoma. A 30-year-old man had a diffuse and poorly defined epigastric mass. Further examination revealed asymmetrical scrotal enlargement. As part of her differential diagnosis, the resident considered the possibility that the man had testicular cancer with regional abdominal para-aortic nodal involvement, the lateral aortic or lumbar nodes. A primary testicular neoplasm is the most common tumor in men between the ages of 25 and 34 and accounts for between 1% and 2% of all malignancies in men. A family history of testicular cancer and maldescent of the testis are strong predisposing factors. Spread of the tumor is typically to the lymph node chains that drain the testes. The testes develop from structures adjacent to the renal vessels in the upper abdomen between the transversalis fascia and the peritoneum. They normally migrate through the inguinal canals into the scrotum just before birth. The testes take with them their arterial supply, their venous drainage, their nerve supply, and their lymphatics. A computed tomography scan revealed a para-aortic lymph node mass in the upper abdomen and enlarged lymph nodes throughout the internal and common iliac lymph node chains. Assuming the scrotal mass was a carcinoma of the testes, which would normally drain into the lateral aortic lumbar nodes in the upper abdomen, it would be very unusual for iliac lymphadenopathy to be present. Further examination of the scrotal mass was required. A transillumination test of the scrotum on the affected side was positive. An ultrasound scan revealed normal right and left testes and a large fluid collection around the right testis. A diagnosis of a right-sided hydrocele was made. Scrotal masses are common in young males, and determining the exact anatomical site of the scrotal mass is of utmost clinical importance. Any mass that arises from the testis should be investigated to exclude testicular cancer. Masses that arise from the epididymis and scrotal lesions such as fluid hydrocele or hernias are also clinically important but are not malignant. The ultrasound scan revealed fluid surrounding the testis, which is diagnostic of a hydrocele. Simple cysts arising from and around the epididymis, epididymal cysts, can be easily defined. A diagnosis of lymphoma was suspected. Lymphoma is a malignant disease of lymph nodes. Most lymphomas are divided into two specific types, namely Hodgkin's lymphoma and non-Hodgkin's lymphoma. If caught early, the prognosis following radical chemotherapy is excellent. The patient underwent a biopsy, which was performed from the posterior approach. He was placed in the prone position in the computed tomography CT scanner. A fine needle with a special cutting device was used to obtain a lymph node sample. A left-sided approach was used because the inferior vena cava is on the right side and the nodes were in the para-aortic regions, i.e., the biopsy needle would have to pass between the inferior vena cava and the aorta from a posterior approach, which is difficult. The skin was anesthetized using local anesthetic at the lateral border of the quadratus lumborum muscle. The needle was angled at approximately 45 dig within the quadratus lumborum muscle and entered the retroperitoneum to lie beside the left-sided para-aortic lymph nodes. Because this procedure is performed using CT guidance, the operator can advance the needle slowly, taking care not to hit other retroperitoneal structures. Good biopsy was obtained, and the diagnosis was Hodgkin's lymphoma. The patient underwent chemotherapy, and 2 years later is in full remission and leads an active life. Case 7. Inguinal hernia. A 35-year-old man had a soft mass approximately 3 cm in diameter in the right scrotum. The diagnosis was a right indirect inguinal hernia. What were the examination findings? The mass was not tender, and the physician was not able to jet above it. The testes were felt separate from the mass, and a transillumination test, in which a bright light is placed behind the scrotum and the scrotal sac is viewed from the front, was negative. A positive test occurs when the light penetrates through the scrotum. When the patient stood up, a positive cough on impulse was felt within the mass. Case 8. Ureteric stone. A 25-year-old man developed severe pain in the left lower quadrant of his abdomen. The pain was diffuse and relatively constant, but did ease for short periods of time. On direct questioning, the patient indicated that the pain was in the inguinal region and radiated posteriorly into his left infrascapular region, loin. A urine dipstick was positive for blood hematuria. A diagnosis of a ureteric stone calculus was made. The patient's initial infrascapular pain, which later radiated to the left groin, relates to passage of the ureteric stone along the ureter. The origin of the pain relates to urethral distension. A series of peristaltic waves along the ureter transport urine along the length of the ureter from the kidney to the bladder. As the ureteric stone obstructs the kidney, the ureter becomes distended, resulting in an exacerbation of the pain. The peristaltic waves are superimposed upon the distension, resulting in periods of exacerbation and periods of relief. The pain is referred. The visceral afferent sensory nerve fibers from the ureter pass into the spinal cord, entering the first and second lumbar segments of the spinal cord. Pain is thus referred to cutaneous regions innervated by somatic sensory nerves from the same spinal cord levels. After careful and delicate maneuvering, the mass could be massaged into the inguinal canal, so emptying from the scrotum. When the massaging hand was removed, the mass recurred in the scrotum. An indirect inguinal hernia enters the inguinal canal through the deep inguinal ring. It passes through the inguinal canal to exit through the superficial inguinal ring in the aponeurosis of the external oblique muscle. The hernia sac lies superior and medial to the pubic tubercle and enters into the scrotum within the spermatic cord. A direct inguinal hernia passes directly through the posterior wall of the inguinal canal. It does not pass down the inguinal canal. If large enough, it may pass through the superficial inguinal ring and into the scrotum. The patient was investigated by a CT scan. Traditionally, a plain radiograph was used to look for the radiopaque stone. 90% of renal stones are radiopaque, and this often proceeded to intravenous urography to determine precise location of renal stones. Currently, low-dose CT of the collecting system is used to visualize the renal stones and pinpoint the level of obstruction using low radiation dose and no intravenous contrast. An ultrasound scan may also be useful to assess for pelvic-calyceal dilation and may reveal stones at the pelviuretral junction or the vesicoureteric junction. Ultrasound is also valuable for assessing other causes of obstruction, e.g., tumors at and around the ureteric orifices in the bladder, and is particularly useful in pregnant women when imaging with the use of radiation is a concern. Usually an intravenous urogram would be carried out to enable assessment of the upper urinary tracts and precise location of the stone. Not infrequently, CT scans of the abdomen are also obtained. These scans not only give information about the kidneys, ureters, and bladder, but also show the position of the stone and other associated pathology. If this patient's infrascapular pain was on the right and predominantly within the right lower abdomen, Appendicitis would also have to be excluded. A CT scan would enable differentiation of appendicitis and urinary colic. Case 9, intra-abdominal abscess. A 27-year-old woman was admitted to the surgical ward with appendicitis. She underwent an appendectomy. It was noted at operation that the appendix had perforated, and there was pus within the abdominal cavity. The appendix was removed and the stump tied. The abdomen was washed out with warm saline solution. The patient initially made an uneventful recovery, but by day 7 she had become unwell, with pain over her right shoulder and spiking temperatures. This patient had developed an intra-abdominal abscess. Any operation on the bowel may involve peritoneal contamination with fecal contents and fecal flora. This may not be appreciated at the time of the operation. Over the postoperative period, an inflammatory reaction ensued and an abscess cavity developed, filling with pus. Typically, the observation chart revealed a swinging pyrexia fever. The most common sites for abscess to develop are the pelvis and the hepatorenal recess. When a patient is in the supine position, the lowest points in the abdominal and pelvic cavities are the posterior superior aspect of the peritoneal cavity, the hepatorenal recess, and in women, the rectouterine pouch of Douglas. The shoulder pain suggested that the abscess was in the hepatorenal recess and that the pain was referred from the diaphragm. The motor and sensory innervation of the diaphragm is from nerves C3 to C5. The somatic pain sensation from the parietal peritoneum covering the undersurface of the diaphragm is carried into the spinal cord by the phrenic nerve C3 to C5 and is interpreted by the brain as coming from skin over the shoulder, a region supplied by other somatic sensory nerves entering the same levels of the spinal cord as those from the diaphragm. A chest radiograph demonstrated elevation of the right hemidiaphragm. This elevation of the right hemidiaphragm was due to the pus tracking from the hepatorenal space around the lateral and anterior aspect of the liver to sit on top of the liver in a subphrenic position. An ultrasound scan demonstrated this collection of fluid. The abscess cavity could be clearly seen by placing the ultrasound probe between ribs G and Schwoll. The inferior border of the right lower lobe lies at rib X in the midmaxillary line. When the probe is placed between ribs G and Schwoll, the ultrasound waves pass between the intercostal muscles and the parietal pleura laterally on the chest wall and continue through the parietal pleura overlying the diaphragm into the cavity of the abscess, which lies below the diaphragm. Drainage was not done by an intercostal route. Instead, using CT guidance and local anesthesia, a subcostal drain was established and 1 liter of pus was removed, EFIG 4.188. It is important to bear in mind that placing a drain through the pleural cavity into the abdominal cavity effectively allows intra-abdominal pus to pass into the thoracic cavity, and that this may produce an empyema of pus in the pleural space. The patient made a slow and uneventful recovery. EFIG 4.188, subphrenic collection of pus and gas, computed tomogram in the axial plane. Case 10. A 45-year-old man developed a low-grade rectal carcinoma just above the anorectal margin. He underwent an abdominoperineal resection of the tumor and was left with a left lower abdominal colostomy, see below. Unfortunately, the man's wife left him for a number of reasons, including lack of sexual desire. He had turned to drink, and over the ensuing years developed cirrhosis. He was brought into the emergency room with severe bleeding from enlarged veins around his colostomy. An emergency transjugular intrahepatic portosystemic shunt was created, which stopped all bleeding EFIGs, 4.189 and 4.190. He is now doing well in a rehabilitation program. A colostomy was necessary because of the loci of the tumor. Carcinoma of the colon and rectum usually develops in older patients, but some people do get tumors early in life. Most tumors develop from benign polyps, which undergo malignant change. As the malignancy develops, it invades through the wall of the bowel and then metastasizes to local lymphatics. The tumor extends within the wall for a few centimeters above and below its origin. Lymphatic spread is to local and regional lymph nodes, and then to the pre-aortic, EFIG, 4.189 position of a transjugular intrahepatic portosystemic shunt stent, radiograph, lymph node chain. These drain eventually into the thoracic duct. When this man was assessed for surgery, the tumor was so close to the anal margin that resection of the sphincters was necessary to be certain that the tumor margins were clear. The bowel cannot be joined to the anus without sphincters because the patient would be fecally incontinent. At surgery, the tumor was excised, including the local regional lymph node chains and the peritumoral fat around the rectum. The free end of the sigmoid colon was brought through a hole in the anterior abdominal wall. The bowel was then carefully sutured to the anterior abdominal wall to allow placement of a bag to collect the feces. This is a colostomy. Contrary to their usual immediate negative reaction to having a bag on the anterior abdominal wall, most patients cope extremely well, especially if they have been cured of cancer. This patient's pelvic nerves were damaged. The radical pelvic surgical dissection damaged the pelvic parasympathetic nerve supply necessary for erection of the penis. Unfortunately, this was not well explained to the patient, which in some part led to the failure of his EFIG, 4.19 functioning transjugular intrahepatic portosystemic shunt, venogram, case 10, Contide, relationship. With any radical surgery in the pelvis, the nerves that supply the penis or clitoris may be damaged, so interfering with sexual function. This patient was bleeding from stomovaresis. As he developed a serious drinking problem, his liver became cirrhotic, and this damaged the normal liver architecture. This in turn increased the blood pressure in the portal vein, portal hypertension. In patients with portal hypertension, small anastomoses develop between the veins of the portal system and the veins of the systemic circulation. These portosystemic anastomoses are usually of little consequence, however. At the gastroesophageal junction, they lie in a submucosal and mucosal position and are subject to trauma. Torrential hemorrhage may occur from even minor trauma, and death may ensue following blood loss. These varices require urgent treatment, which includes injecting sclerosant substances, banding, and even surgical ligation. Fortunately, most of the other portosystemic anastomoses are of relatively little consequence. In patients with colostomies, small veins may develop between the veins of the large bowel portal system drainage and cutaneous veins on the anterior abdominal wall systemic veins. If these veins become enlarged because of portal hypertension, they are subject to trauma as feces are passed through the colostomy. Torrential hemorrhage may ensue if they are damaged. Case 11, caval obstruction. A 62-year-old man came to the emergency department with swelling of both legs and a large left varicocele, enlarged and engorged varicose veins around the left testis and within the left pampiniform plexus of veins. The patient was known to have a left renal cell carcinoma and was due to have this operated on the following week. Anatomically, it is possible to link all of the findings with the renal cell carcinoma by knowing the biology of the tumor. Renal cell carcinoma tends to grow steadily and predictably. Typically, when the tumor is less than 3 to 4 cm, it remains confined to the kidney. Large tumors have the propensity to grow into the renal vein, the inferior vena cava, and the right atrium, and through the heart into the pulmonary artery. The tumor grew into the renal vein. As the tumor grew into the renal vein, it blocked off all tributaries draining into the vein, the largest of which is a procedure was carried out to lower the portal pressure. To reduce the pressure in the portal vein in this patient, several surgical procedures were considered. These included sewing the side of the portal vein onto the inferior vena cava portacaval shunt, and sewing the splenic vein onto the renal vein, a splenorenal shunt. These procedures, however, require a large abdominal incision and are extremely complex. As an alternative, it was decided to create a transjugular intrahepatic portosystemic shunt. Creating a transjugular intrahepatic portosystemic shunt is a relatively new technique that may be carried out under local anesthesia. Using a right internal jugular approach, a long needle is placed through the internal jugular vein, the superior vena cava, and the right atrium into the inferior vena cava. The right hepatic vein is cannulated, and with special steering wires, a needle is passed through the hepatic substance directly into the right branch of the portal vein. A small balloon is passed over the wire and through the hepatic substance and is inflated. After the balloon has been removed, a metallic stent, a flexible wire tube, is placed across this tract in the liver to keep it open. Blood now freely flows from the portal vein into the right hepatic vein, creating a portal systemic shunt. As a result of this procedure, the pressure in this patient's portal system is lower and similar to that of the systemic venous system, so reducing the potential for bleeding at the portosystemic anastomosis, i.e. the colostomy, left testicular vein. This blockage of the left testicular vein caused a dilation of the veins around the left testis. A varicose cell occurred. The swollen legs were accounted for by caval obstruction. The tumor grew along the renal vein and into the inferior vena cava toward the heart. Renal tumors can grow rapidly. In this case, the tumor grew rapidly into the inferior vena cava, occluding it. This increased the pressure in the leg veins, resulting in swelling and pitting edema of the ankles. The patient unfortunately died on the operating table. In this patient's case, a tongue of tumor grew into the inferior vena cava. At the time of surgery, the initial dissection mobilized the kidney on its vascular pedicle. However, a large portion of tumor became detached in the inferior vena cava. The tumor embolus passed through the right atrium and right ventricle and occluded the pulmonary artery. This could not be cleared at the time of surgery, and the patient succumbed. Case 12, diverticular disease. A 65-year-old businessman came to the emergency department with severe lower abdominal pain that was predominantly central and left-sided. He had pain radiating into the left loin, and he also noticed he was passing gas and fecal debris as he urinated. A CT scan of his abdomen and pelvis was performed, EFIG 4191. The CT scan demonstrated a collection of fluid, likely a pelvic abscess in the left iliac fossa. Associated with this collection of fluid was significant bowel wall thickening of the sigmoid colon and multiple small diverticula arising throughout the sigmoid colon. Gas was present in the bladder. An obstruction was noted in the left ureter and the left pelvic lysal system. The patient underwent an urgent operation as the surgeons entered into the abdominal cavity through a midline incision. The tissues in the left iliac fossa were EFIG 4.191. A computed tomogram in the axial plane of the pelvis demonstrates a loop of sigmoid colon with numerous diverticula and a large abscess in the pelvic cavity, significantly inflamed. The surgeon used his hand to mobilize the sigmoid colon and entered a cavity from which there was a whoosh of pus, as indicated on the CT scan. The pus was washed out and drained. The sigmoid colon was remarkably thickened and inflamed and stuck to the dome of the bladder. Careful finger dissection revealed a small perforation in the dome of the bladder, allowing the passage of fecal material and gas into the bladder and producing the patient's symptoms of pneumaturia and fecaluria. The sigmoid colon was resected. The rectal stump was oversewn, and the descending colon was passed through the anterior abdominal wall to form a colostomy. The bladder was catheterized, and the small hole in the dome of the bladder was oversewn. The patient had a difficult postoperative period in the intensive care unit where he remained parectual and septic. The colostomy began to function well. An ultrasound was performed and demonstrated the continued dilation in the left kidney, and the patient underwent a nephrostomy. Under ultrasound guidance, a drainage catheter was placed into the renal pelvis through the renal cortex on the left. A significant amount of pus was drained from the renal tract initially, however. After 24 hours, urine passed freely. The likely cause for the obstruction was the inflammation around the distal ureter on the left. It is also possible that a small ureteric perforation occurred, allowing bacteria to enter the urinary tract. The patient made a further uneventful recovery with resumption of normal renal function and left the hospital. On return to the surgeon in the outpatient clinic some weeks later, the patient did not wish to continue with his colostomy and bag. Further to discussion, Surgery was planned to join the patient. At operation, the colostomy was taken down, and the rectal stump was identified. There was, however, a significant gap between the bowel ends. To enable the bowel to be sutured, the descending colon was mobilized from the posterior abdominal wall. An anastomosis was performed, and the patient left the hospital 1 week later and currently remains well. Case 13. Endoleak after endovascular repair of abdominal aortic aneurysm. A 72-year-old man was brought to the emergency department with an abdominal aortic aneurysm, an expansion of the infrarenal abdominal aorta. The aneurysm measured 10 cm, and after discussion with the patient, it was scheduled for repair. The surgical and endovascular treatment options were explained to the patient. Treatment of abdominal aortic aneurysms has been for many years an operative procedure where the dilation ballooning of the aorta is resected and a graft is sewn into position. A modern option is to place a graft to line the aneurysm from within the artery. Endovascular aneurysm repair. In this technique, the surgeon dissects the femoral artery and makes a small hole in it. The graft is compressed within a catheter, and the catheter is passed through the femoral artery and the iliac arterial system into the distal abdominal aorta. The graft can then be released inside the aorta, effectively relining it to prevent further expansion of the aneurysm. Occasionally, the relined aneurysm may continue to enlarge after the endovascular graft has been placed and a cause needs to be identified. A Doppler ultrasound investigation of the abdomen and a CT scan revealed there was flow between the endovascular lining and the wall of the aneurysm. The likely sources for this bleeding were assessed. The graft usually begins below the level of the renal arteries and divides into 2 limbs that end in the common iliac arteries. The aneurysm may continue to be fed from any vessels between the graft and the aneurysm wall. These vessels can include the lumbar arteries and the inferior mesenteric artery. Interestingly, blood usually flows from the abdominal aorta into the inferior mesenteric artery and the lumbar arteries. However, with the changes in flow dynamics with the graft in place, blood may flow in the opposite direction through these branches, thereby leading to enlargement of the aneurysm. Blood flow was from the superior mesenteric artery into the aneurysm sac. Above the level of the graft, the superior mesenteric artery arises normally. From the right colic and middle colic branches, a marginal branch around the colon anastomoses in the region of the splenic flexure, with marginal branches from the inferior mesenteric artery. This can become a hypertrophied vessel known as the marginal artery of Drummond. In this situation, blood passed retrogradely into the inferior mesenteric artery, filling the aneurysm and allowing it to remain pressurized and expand. The inferior mesenteric artery was ligated laparoscopically, and the aneurysm failed to expand further. Over the ensuing 6 months, the aneurysm contracted. The patient remains fit and healthy with 2 small scars in the groin. Conceptual overview, general description. The pelvis and perineum are interrelated regions associated with the pelvic bones and terminal parts of the vertebral column. The pelvis is divided into 2 regions. In the superior region related to upper parts of the pelvic bones and lower lumbar vertebrae is the false pelvis, greater pelvis, and is generally considered part of the abdominal cavity fig. 5.1. The true pelvis, lesser pelvis, is related to the inferior parts of the pelvic bones, sacrum coccyx, and has an inlet and an outlet. The bowl-shaped pelvic cavity enclosed by the true pelvis consists of the pelvic inlet, walls, and floor. This cavity is continuous superiorly with the abdominal cavity and contains elements of the urinary, gastrointestinal, and reproductive systems. The perineum fig 5.1 is inferior to the floor of the pelvic cavity. Its boundaries form the pelvic outlet. The perineum contains the external genitalia and external openings of the genitourinary and gastrointestinal systems. Functions: contains and supports the bladder, rectum, anal canal, and reproductive tracts. Within the pelvic cavity, the bladder is positioned anteriorly and the rectum posteriorly in the midline, As it fills, the bladder expands superiorly into the abdomen. It is supported by adjacent elements of the pelvic bone and by the pelvic floor. The urethra passes through the pelvic floor to the perineum, where in women it opens externally Fig 5.2a, and in men it enters the base of the penis, Fig 5.2b. Continuous with the sigmoid colon at the level of vertebra CA, the rectum terminates at the anal canal, which penetrates the pelvic floor to open into the perineum. The anal canal is angled posteriorly on the rectum. This flexure is maintained by muscles of the pelvic floor and is relaxed during defecation. A skeletal muscle sphincter is associated with the anal canal and the urethra as each passes through the pelvic floor. The pelvic cavity contains most of the reproductive tract in women and part of the reproductive tract in men. In women, the vagina penetrates the pelvic floor and connects with the uterus in the pelvic cavity. The uterus is positioned between the rectum and the bladder. A uterine fallopian tube extends laterally on each side toward the pelvic wall to open near the ovary. In men, the pelvic cavity contains the site of connection between the urinary and reproductive tracts. It also contains major glands associated with the reproductive system, the prostate, and 2 seminal vesicles, Figure 5.2. The pelvis and perineum contain and support terminal parts of the gastrointestinal, urinary, and reproductive systems. A. In women, 416 billions. In men, anchors the roots of the external genitalia. In both genders, the roots of the external genitalia, the clitoris, and the penis are firmly anchored to a bony margin of the anterior half of the pelvic outlet and a thick fibrous perineal membrane, which fills the area. Fig 5.3. The roots of the external genitalia consist of erectile vascular tissues and associated skeletal muscles. Component parts. Pelvic inlet. The pelvic inlet is somewhat heart-shaped and completely ringed by bone. Fig 5.4. Posteriorly, the inlet is bordered by the body of vertebrae, which projects into the inlet as the sacral promontory. On each side of this vertebra, wing-like transverse processes called the alae wings contribute to the margin of the pelvic inlet. Laterally, a prominent rim on the pelvic bone continues the boundary of the inlet forward to the pubic symphysis, where the 2 pelvic bones are joined in the midline. Structures pass between the pelvic cavity and the abdomen through the pelvic inlet. During childbirth, the fetus passes through the pelvic inlet from the abdomen, into which the uterus has expanded during pregnancy, and then passes through the pelvic outlet, pelvic walls. The walls of the true pelvis consist predominantly of bone, muscle, and ligaments, with the sacrum, coccyx, and inferior half of the pelvic bones forming much of them. 2 ligaments, the sacrospinous and the sacrotuberous ligaments, are important architectural elements of the walls because they link each pelvic bone to the sacrum and coccyx, Figure 5.5a. These ligaments also convert 2 notches on the pelvic bones, the greater and lesser sciatic notches, into foramina on the lateral pelvic walls. Completing the walls are the obturator, internus, and piriformis muscles, Figure 5.5b, which arise in the pelvis and exit through the sciatic foramina to act on the hip joint, Figure 5.5, pelvic walls. A. Bones and ligaments of the pelvic walls. B. Muscles of the pelvic walls, pelvic outlet. The diamond-shaped pelvic outlet is formed by both bone and ligaments, Figure 5.6. It is limited anteriorly in the midline by the pubic symphysis. On each side, the inferior margin of the pelvic bone projects posteriorly and laterally from the pubic symphysis to end in a prominent tuberosity, the ischial tuberosity. Together, these elements construct the pubic arch, which forms the margin of the anterior half of the pelvic outlet. The sacrotuberous ligament continues this margin posteriorly from the ischial tuberosity to the coccyx and sacrum. The pubic symphysis, ischial tuberosities, and coccyx can all be palpated. Pelvic floor. The pelvic floor, which separates the pelvic cavity from the perineum, is formed by muscles and fascia. Fig 5.7, Two levator ani muscles attach peripherally to the pelvic walls and join each other at the midline by a connective tissue raphe. Together, they are the largest components of the bowl or funnel-shaped structure known as the pelvic diaphragm, which is completed posteriorly by the coccygeus muscles. These latter muscles overlie the sacrospinous ligaments and pass between the margins of the sacrum and the coccyx and a prominent spine on the pelvic bone, the ischial spine. The pelvic diaphragm forms most of the pelvic floor and in its anterior regions contains a U-shaped defect which is associated with elements of the urogenital system. The anal canal passes from the pelvis to the perineum through a posterior circular orifice in the pelvic diaphragm. The pelvic floor is supported anteriorly by the perineal membrane and in muscles in the deep perineal pouch. The perineal membrane is a thick triangular fascial sheet that fills the space between the arms of the pubic arch and has a free posterior border, Fig 5.7. The deep perineal pouch is a narrow region superior to the perineal membrane. The margins of the U-shaped defect in the pelvic diaphragm merge into the walls of the associated viscera and with muscles in the deep perineal pouch below. The vagina and the urethra penetrate the pelvic floor to pass from the pelvic cavity to the perineum. Pelvic cavity. The pelvic cavity is lined by peritoneum continuous with the perineum of the abdominal cavity that drapes over the superior aspects of the pelvic viscera, but in most regions does not reach the pelvic floor, figure 5.8a. The pelvic viscera are located in the midline of the pelvic cavity. The bladder is anterior and the rectum is posterior. In women, the uterus lies between the bladder and rectum, figure 5.8b. Other structures, such as vessels and nerves, lie deep to the peritoneum in association with the pelvic walls and on either side of the pelvic viscera, figure 5.8 pelvic cavity and peritoneum. A in men, sagittal section. B in women, anterior view, perineum. The perineum lies inferior to the pelvic floor between the lower limbs, figure 5.9. Its margin is formed by the pelvic outlet. An imaginary line between the ischial tuberosities divides the perineum into two triangular regions. Anteriorly, the urogenital triangle contains the roots of the external genitalia, and in women, the openings of the urethra and the vagina, fig 5.9a. In men, the distal part of the urethra is enclosed by erectile tissues and opens at the end of the penis, figure 5.9b. Posteriorly, the anal triangle contains the anal aperture. Relationship to other regions. Abdomen. The cavity of the true pelvis is continuous with the abdominal cavity at the pelvic inlet, figure 5.1a. All structures passing between the pelvic cavity and abdomen, including major vessels, nerves, and lymphatics, as well as the sigmoid colon and ureters pass via the inlet. In men, the ductus deferens on each side passes through the anterior abdominal wall and over the inlet to enter the pelvic cavity. In women, ovarian vessels, nerves, and lymphatics pass through the inlet to reach the ovaries, which lie on each side just inferior to the pelvic inlet. Figure 5.10 areas of communication between the true pelvis and other regions. A. Between the true pelvis, abdomen, and lower limb. Lower limb, 3 apertures in the pelvic wall communicate with the lower limb. Figure 5.10a. An obturator canal, the greater sciatic foramen, and the lesser sciatic foramen. The obturator canal forms a passageway between the pelvic cavity and the adductor region of the thigh and is formed in the superior aspect of the obturator foramen. The lesser sciatic foramen formed in the superior aspect of the obturator. 3 apertures in the pelvic wall communicate with the lower limb. Figure 5.10a, the obturator canal, the greater sciatic foramen, and the lesser sciatic foramen. The obturator canal forms a passageway between the pelvic cavity and the adductor region of the thigh, and is formed in the superior aspect of the obturator foramen, between bone, a connective tissue membrane, and muscles that fill the foramen. The lesser sciatic foramen, which lies inferior to the pelvic floor, provides communication between the gluteal region and the perineum, figure 5.10b. The pelvic cavity also communicates directly with the perineum through a small gap between the pubic symphysis and the perineal membrane, fig 510b. Key features: the pelvic cavity projects posteriorly. In the anatomical position, the anterior superior iliac spines and the superior edge of the pubic symphysis lie in the same vertical plane, figure 5.11. Consequently, the pelvic inlet is angled 50 degrees 60 degree forward relative to the horizontal plane, and the pelvic cavity projects posteriorly from the abdominal cavity. Meanwhile, the urogenital part of the pelvic outlet, the pubic arch, is oriented in a nearly horizontal plane, whereas the posterior part of the outlet is positioned more vertically. The urogenital triangle of the perineum therefore faces inferiorly, while the anal triangle faces more posteriorly. Figure 5.1, orientation of the pelvis and pelvic cavity in the anatomical. Important structures cross the ureters in the pelvic cavity. The ureters drain the kidneys, course down the posterior abdominal wall, and cross the pelvic inlet to enter the pelvic cavity. They continue inferiorly along the lateral pelvic wall and ultimately connect with the base of the bladder. An important structure crosses the ureters in the pelvic cavity in both men and women. In women, the uterine artery crosses the ureter lateral to the cervix of the uterus, figure 512a, and in men, the ductus deferens crosses over the ureter just posterior to the bladder, figure 512b. The prostate in men and the uterus in women are anterior to the rectum. In men, the prostate gland is situated immediately anterior to the rectum, just above the pelvic floor, figure 513. It can be felt by digital palpation during a rectal examination. In both sexes, the anal canal and the lower rectum also can be evaluated during a rectal examination by a clinician. In women, the cervix and lower part of the body of the uterus also are palpable. However, these structures can more easily be palpated with a bimanual examination, where the index and middle fingers of a clinician's hand are placed in the vagina and the other hand is placed on the lower anterior abdominal wall. The organs are felt between the two hands. This bimanual technique can also be used to examine the ovaries and uterine tubes. The perineum is innervated by sacral spinal cord segments. Dermatomes of the perineum in both men and women are from spinal cord levels S3 to S5, except for the anterior regions, which tend to be innervated by spinal cord level L1 by nerves associated with the abdominal wall, figure 5.4. Dermatomes of L2 to S2 are predominantly in the lower limb. Most of the skeletal muscles contained in the perineum and the pelvic floor, including the external anal sphincter and external urethral sphincter, are innervated by spinal cord levels S2 to S4. Much of the somatic motor and sensory innervation of the perineum is provided by the pudendal nerve from spinal cord levels S2 to S4. Nerves are related to bone. The pudendal nerve is the major nerve of the perineum and is directly associated with the ischial spine of the pelvis, figure 5.15. On each side of the body, these spines and the attached sacrospinous ligaments separate the greater sciatic foramina from the lesser sciatic foramina on the lateral pelvic wall. The pudendal nerve leaves the pelvic cavity through the greater sciatic foramen and then immediately enters the perineum inferiorly to the pelvic floor by passing around the ischial spine and through the lesser sciatic foramen, figure 5.15. The ischial spine can be palpated transvaginally in women and is the landmark that can be used for administering a pudendal nerve block. Parasympathetic innervation from spinal cord levels S2 to S4 controls erection. The parasympathetic innervation from spinal cord levels 2 to S4 controls genital erection in both women and men. Figure 516. On each side, preganglionic parasympathetic nerves leave the anterior rami of the sacrospinal nerves and enter the inferior hypogastric plexus pelvic plexus on the lateral pelvic wall. The two inferior hypogastric plexuses are inferior extensions of the abdominal prevertebral plexus that forms on the posterior abdominal wall in association with the abdominal aorta. Nerves derived from these plexuses penetrate the pelvic floor to innervate the erectile tissues of the clitoris in women and the penis in men. Muscles and fascia of the pelvic floor and perineum intersect at the perineal body. Structures of the pelvic floor intersect with structures in the perineum at the perineal body, figure 5.17. This poorly defined fibromuscular node lies at the center of the perineum, approximately midway between the two ischial tuberosities. Converging at the perineal body are 1. The levator ani muscles of the pelvic diaphragm, and muscles in the urogenital and anal triangles of the perineum, including the skeletal muscle sphincters associated with the urethra, vagina, and anus. The course of the urethra is different in men and women. In women, the urethra is short and passes inferiorly from the bladder through the pelvic floor and opens directly into the perineum, figure 5.18a. In men, the urethra passes through the prostate before coursing through the deep perineal pouch and perineal membrane, and then becomes enclosed within the erectile tissues of the penis before opening at the end of the penis, figure 5.18b. The penile part of the male urethra has two angles. The more important of these is a fixed angle where the urethra bends anteriorly in the root of the penis after passing through the perineal membrane. Another angle occurs distally where the unattached part of the penis curves inferiorly. When the penis is erect, this second angle disappears. It is important to consider the different courses of the urethra in men and women when catheterizing patients and when evaluating perineal injuries and pelvic pathology. Regional anatomy. The pelvis is the region of the body surrounded by the pelvic bones and the inferior elements of the vertebral column. It is divided into two major regions. The superior region is the false greater pelvis and is part of the abdominal cavity. The inferior region is the true lesser pelvis, which encloses the pelvic cavity. The bowl-shaped pelvic cavity is continuous above with the abdominal cavity. The rim of the pelvic cavity, the pelvic inlet, is completely encircled by bone. The pelvic floor is a fibromuscular structure separating the pelvic cavity above from the perineum below. The perineum is inferior to the pelvic floor, and its margin is formed by the pelvic outlet. The perineum contains the terminal openings of the gastrointestinal and urinary systems, the external opening of the reproductive tract, and the roots of the external genitalia. Pelvis, bones. The bones of the pelvis consist of the right and left pelvic hip bones, the sacrum, and the coccyx. The sacrum articulates superiorly with vertebra LV at the lumbosacral joint. The pelvic bones articulate posteriorly with the sacrum at the sacroiliac joints, and with each other anteriorly at the pubic symphysis. Pelvic bone. The pelvic bone is irregular in shape and has two major parts separated by an oblique line on the medial surface of the bone, figure 5.19a. The pelvic bone above this line represents the lateral wall of the false pelvis, which is part of the abdominal cavity. The pelvic bone below this line represents the lateral wall of the true pelvis, which contains the pelvic cavity. The linea terminalis is the lower 2/3 of this line and contributes to the margin of the pelvic inlet. The lateral surface of the pelvic bone has a large articular socket, the acetabulum, which together with the head of the femur forms the hip joint, figure 5.19b. Inferior to the acetabulum is the large obturator foramen, most of which is closed by a flat connective tissue membrane, the obturator membrane. A small obturator canal remains open superiorly between the membrane and adjacent bone, providing a route of communication between the lower limb and the pelvic cavity. The posterior margin of the bone is marked by two notches separated by the ischial spine, and the greater sciatic notch and the lesser sciatic notch. The posterior margin terminates inferiorly as the large ischial tuberosity. The irregular anterior margin of the pelvic bone is marked by the anterior superior iliac spine, the anterior inferior iliac spine, and the pubic tubercle. Components of the pelvic bone. Each pelvic bone is formed by three elements: the ilium, pubis, and ischium. At birth, These bones are connected by cartilage in the area of the acetabulum. Later, at between 16 and 18 years of age, they fuse into a single bone, figure 5.20, ilium. Of the three components of the pelvic bone, the ilium is the most superior in position. The ilium is separated into upper and lower parts by a ridge on the medial surface, figure 5.21a. Posteriorly, the ridge is sharp and lies immediately superior to the surface of the bone that articulates with the sacrum. This sacral surface has a large L-shaped facet for articulating with the sacrum and an expanded posterior roughened area for the attachment of the strong ligaments that support the sacroiliac joint, figure 5.21. Anteriorly, the ridge separating the upper and lower parts of the ilium is rounded and termed the arcuate line. Figure 5.21 components of the pelvic bone: A. Medial surface. B. Lateral surface. The arcuate line forms part of the linea terminalis in the pelvic brim. The portion of the ilium lying inferiorly to the arcuate line is the pelvic part of the ilium and contributes to the wall of the lesser or true pelvis. The upper part of the ilium expands to form a flat fan-shaped wing, which provides bony support for the lower abdomen or false pelvis. This part of the ilium provides attachment for muscles functionally associated with the lower limb. The anteromedial surface of the wing is concave and forms the iliac fossa. The external gluteal surface of the wing is marked by lines and roughenings and is related to the gluteal region of the lower limb, figure 5.21b. The entire superior margin of the ilium is thickened to form a prominent crest, the iliac crest, which is the site of attachment for muscles and fascia of the abdomen, back, and lower limb, and terminates anteriorly as the anterior superior iliac spine and posteriorly as the posterior superior iliac spine. A prominent tubercle, the tuberculum of the iliac crest, projects laterally near the anterior end of the crest. The posterior end of the crest thickens to form the iliac tuberosity. Inferior to the anterior superior iliac spine of the crest, on the anterior margin of the ilium, is a rounded protuberance called the anterior inferior iliac spine. This structure serves as the point of attachment for the rectus femoris muscle of the anterior compartment of the thigh and the iliofemoral ligament associated with the hip joint. A less prominent posterior inferior iliac spine occurs along the posterior border of the sacral surface of the ilium, where the bone angles forward to form the superior margin of the greater sciatic notch. In the clinic, bone marrow biopsy. In certain diseases, e.g. leukemia, a sample of bone marrow must be obtained to assess the stage and severity of the problem. The iliac crest is often used for such bone marrow biopsies. The iliac crest lies close to the surface and is easily palpated. A bone marrow biopsy is performed by injecting anesthetic in the skin and passing a cutting needle through the cortical bone of the iliac crest. The bone marrow is aspirated and viewed under a microscope. Samples of cortical bone can also be obtained in this way to provide information about bone metabolism. Pubis, the anterior and inferior part of the pelvic bone, is the pubis, figure 5.21. It has a body and two arms, rami. The body is flattened dorsoventrally and articulates with the body of the pubic bone on the other side at the pubic symphysis. The body has a rounded pubic crest on its superior surface that ends laterally as the prominent pubic tubercle. The superior pubic ramus projects posterolaterally from the body and joins with the ilium and ischium at its base, which is positioned toward the acetabulum. The sharp superior margin of this triangular surface is termed the pecten pubis pectineal line, which forms part of the linea terminalis of the pelvic bone and the pelvic inlet. Anteriorly, this line is continuous with the pubic crest, which also is part of the linea terminalis and pelvic inlet. The superior pubic ramus is marked on its inferior surface by the obturator groove, which forms the upper margin of the obturator canal. The inferior ramus projects laterally and inferiorly to join with the ramus of the ischium. Ischium. The ischium is the posterior and inferior part of the pelvic bone, figure 5.21. It has a large body that projects superiorly to join with the ilium and the superior ramus of the pubis, and a ramus that projects and anteriorly to join with the inferior ramus of the pubis. Posterior margin of the bone is marked by a prominent ischial spine that separates the lesser sciatic notch below from the greater sciatic notch above. The most prominent feature of the ischium is a large tuberosity. The ischial tuberosity on the posterior-inferior aspect of the bone. This tuberosity is an important site for the attachment of lower limb muscles and for supporting the body when sitting. Sacrum. The sacrum, which has the appearance of an inverted triangle, is formed by the fusion of the 5 sacral vertebrae, figure 5.22. The base of the sacrum articulates with vertebra LV, and its apex articulates with the coccyx. Each of the lateral surfaces of the bone bears a large L-shaped facet for articulation with the ilium of the pelvic bone. Posterior to the facet is a large roughened area for the attachment of ligaments that support the sacroiliac joint. The superior surface of the sacrum is characterized by the superior aspect of the body of vertebrae and is flanked on each side by an expanded wing-like transverse process termed the ALA. The anterior edge of the vertebral body projects forward as the promontory. The anterior surface of the sacrum is concave. The posterior surface is convex. Because the transverse processes of adjacent sacral vertebrae fuse lateral to the position of the intervertebral foramina and lateral to the bifurcation of spinal nerves into posterior and anterior rami. The posterior and anterior rami of spinal nerves, S1 to S4, emerge from the sacrum through separate foramina. There are 4 pairs of anterior sacral foramina on the anterior surface of the sacrum for anterior rami, and 4 pairs of posterior sacral foramina on the posterior surface for the posterior rami. The sacral canal is a continuation of the vertebral canal that terminates as the sacral hiatus, coccyx. The small terminal part of the vertebral column is the coccyx, which consists of 4 fused coccygeal vertebrae, figure 5.22, and, like the sacrum, has the shape of an inverted triangle. The base of the coccyx is directed superiorly. The superior surface bears a facet for articulation with the sacrum and 2 horns, or cornua, 1 on each side, that project upward to articulate or fuse with similar downward projecting cornua from the sacrum. These processes are modified superior and inferior articular processes that are present on other vertebrae. Each lateral surface of the coccyx has a small rudimentary transverse process extending from the first coccygeal vertebra. Vertebral arches are absent from coccygeal vertebrae, therefore no bony vertebral canal is present in the coccyx. In the clinic, pelvic fracture. The pelvis can be viewed as a series of anatomical rings. There are 3 bony rings and 4 fibro-osseous rings. The major bony pelvic ring consists of parts of the sacrum, ilium, and pubis, which forms the pelvic inlet. 2 smaller subsidiary rings are the obturator foramina, the greater and lesser sciatic foramina formed by the greater and lesser sciatic notches, and the sacrospinous and sacrotuberous ligaments form the 4 fibro-osseous rings. The rings, which are predominantly bony, i.e. the pelvic inlet and the obturator foramina, are brittle rings. It is not possible to break one side of the ring without breaking the other side of the ring, which in clinical terms means that if a fracture is demonstrated on one side, a second fracture should always be suspected. Fractures of the pelvis may occur in isolation, however. They usually occur in trauma patients and warrant special mention. Owing to the large bony surfaces of the pelvis, a fracture produces an area of bone that can bleed significantly. A large hematoma may be produced, which can compress organs such as the bladder and the ureters. This blood loss may occur rapidly, reducing the circulating blood volume, and, unless this is replaced, the patient will become hypovolemic and shock will develop. Pelvic fractures may also disrupt the contents of the pelvis, leading to urethral disruption, potential bowel rupture, and nerve damage. Joints, lumbosacral joints. The sacrum articulates superiorly with the lumbar part of the vertebral column. The lumbosacral joints are formed between vertebra LV and the sacrum and consist of the two zygapophyseal joints, which occur between adjacent inferior and superior articular processes, and an intervertebral disc that joins the bodies of vertebrae LV and psi, figure 5.23a. These joints are similar to those between other vertebrae, with the exception that the sacrum is angled posteriorly on vertebra LV. As a result, the anterior part of the intervertebral disc between the two bones is thicker than the posterior part. The lumbosacral joints are reinforced by strong iliolumbar and lumbosacral ligaments that extend from the expanded transverse processes of vertebra LV to the ilium and the sacrum, respectively, figure 5.23b. Sacroiliac joints. The sacroiliac joints transmit forces from the lower limbs to the vertebral column. They are synovial joints between the L-shaped articular facets on the lateral surfaces of the sacrum and similar facets on the iliac parts of the pelvic bones, figure 5.24a. The joint surfaces have an irregular contour and interlock to resist movement. The joints often. Figure 5.24 sacroiliac joints and associated ligaments. A. Lateral view. B. Anterior view. C. Posterior view. Become fibrous with age and may become completely ossified. Each sacroiliac joint is stabilized by three ligaments. The anterior sacroiliac ligament, which is a thickening of the fibrous membrane of the joint capsule, and runs anteriorly and inferiorly to the joint fig 524b. The interosseous sacroiliac ligament, which is the largest, strongest ligament of the three and is positioned immediately posterior-superior to the joint and attaches to adjacent expansive roughened areas on the ilium and sacrum, thereby filling the gap between the two bones, figure 5.24ac, and the posterior sacroiliac ligament, which covers the interosseous sacroiliac ligament, figure 5.24c. Pubic symphysis joint. The pubic symphysis lies anteriorly between the adjacent surfaces of the pubic bones, figure 5.25. Each of the joint surfaces is covered by hyaline cartilage and is linked across the midline to adjacent surfaces by fibrocartilage. The joint is surrounded by interwoven layers of collagen fibers, and the two major ligaments associated with it are the superior pubic ligament located above the joint and the inferior pubic ligament located below it. In the clinic, common problems with the sacroiliac joints. As with many weight-bearing joints, degenerative changes may occur with the sacroiliac joints and cause pain and discomfort in the region. In addition, disorders associated with the major histocompatibility complex antigen HLA-B27, such as ankylosing spondylitis, psoriatic arthritis, inflammatory arthritis, associated with inflammatory bowel disease and reactive arthritis, the group referred to as seronegative spondyloarthropathies, can produce specific inflammatory changes within these joints. Orientation. In the anatomical position, the pelvis is oriented so that the front edge of the top of the pubic symphysis and the anterior superior iliac spines lie in the same vertical plane, figure 5.26. As a consequence, the pelvic inlet, which marks the entrance to the pelvic cavity, is tilted to face anteriorly, and the bodies of the pubic bones and the pubic arch are positioned in a nearly horizontal plane facing the ground. Differences between men and women. The pelvises of women and men differ in a number of ways, many of which have to do with the passing of a baby through a woman's pelvic cavity during childbirth. The pelvic inlet in women is circular, figure 5.27a, compared with the heart-shaped pelvic inlet, figure 5.27b in men. The more circular shape is partly caused by the less distinct promontory and broader alae in women. The angle formed by the two arms of the pubic arch is larger in women, 80 degree, 85 degree, than it is in men, 50 degree, 60 degree. The ischial spines generally do not project as far medially into the pelvic cavity in women as they do in men. Men, figure 5.2, 7 structure of the bony pelvis. A. In women. B. In men. The angle formed by the pubic arch can be approximated by the angle between the thumb and index finger for women, and the angle between the index finger and middle finger for men, as shown in the insets. True pelvis. The true pelvis is cylindrical and has an inlet, a wall, and an outlet. The inlet is open, whereas the pelvic floor closes the outlet and separates the pelvic cavity above from the perineum below. Pelvic inlet. The pelvic inlet is the circular opening between the abdominal cavity and the pelvic cavity through which structures traverse between the abdomen and pelvic cavity. It is completely surrounded by bones and joints. Figure 5.28. The promontory of the sacrum protrudes into the inlet, forming its posterior margin in the midline. On either side of the promontory, the margin is formed by the alley of the sacrum. The margin of the pelvic inlet then crosses the sacroiliac joint and continues along the linea terminalis, i.e. the arcuate line, the pecten pubis or pectineal line, and the pubic crest to the pubic symphysis. Pelvic wall. The walls of the pelvic cavity consist of the sacrum, the coccyx, the pelvic bones inferior to the linea terminalis, 2 ligaments and 2 muscles, ligaments of the pelvic wall. The sacrospinous and sacrotuberous ligaments, figure 5.29a, are major components of the lateral pelvic walls that help define the apertures between the pelvic cavity and adjacent regions through which structures pass. The smaller of the two, the sacrospinous ligament, is triangular, with its apex attached to the ischial spine and its base attached to the related margins of the sacrum and the coccyx. The sacrotuberous ligament is also triangular and is superficial to the sacrospinous ligament. Its base has a broad attachment that extends from the posterior superior iliac spine of the pelvic bone, along the dorsal aspect and the lateral margin of the sacrum, and onto the dorsolateral surface of the coccyx. Laterally, the apex of the ligament is attached to the medial margin of the ischial tuberosity. These ligaments stabilize the sacrum on the pelvic bones by resisting the upward tilting of the inferior aspect of the sacrum, figure 5.29b. They also convert the greater and lesser sciatic notches of the pelvic bone into foramina, figure 5.29ab. The greater sciatic foramen lies superior to the sacrospinous ligament and the ischial spine. The lesser sciatic foramen lies inferior to the ischial spine and sacrospinous ligament between the sacrospinous and sacrotuberous ligaments. Muscles of the pelvic wall, 2 muscles, the obturator internus and the piriformis, contribute to the lateral walls of the pelvic cavity. These muscles originate in the pelvic cavity, but attach peripherally to the femur. Obturator internus. The obturator internus is a flat, fan-shaped muscle that originates from the deep surface of the obturator membrane and from associated regions of the pelvic bone that surround the obturator foramen, figure 5.30 in table 5.1, figure 5.2. 9 sacrospinous and sacrotuberous ligaments. A. Medial view of right side of pelvis. B. Function of the ligaments, 442. Fig. 530 obturator internus and piriformis muscles, medial view of right side of pelvis. Table 5.1 muscle obturator internus piriformis muscles of the pelvic walls. Anterolateral wall of true pelvis, deep surface of obturator membrane and surrounding bone, anterior surface of sacrum. Between anterior sacral foraminate insertion, medial surface of greater trochanter, femur medial side, of superior border of greater trochanter, of femur innervation nerve to obturator internus L5, side branches from SI and S2 function lateral, rotation of the extended hip joint, abduction of flexed hip, lateral rotation of the extended hip joint, abduction of flexed hip. The muscle fibers of the obturator internus converge to form a tendon that leaves the pelvic cavity through the lesser sciatic foramen, makes a 90-degree bend, around the ischium between the ischial spine and ischial tuberosity, and then passes posterior to the hip joint to insert on the greater trochanter of the femur. The obturator internus forms a large part of the anterolateral wall of the pelvic cavity, piriformis. The piriformis is triangular and originates in the bridges of bone between the four anterior sacral foramina. It passes laterally through the greater sciatic foramen, crosses the posterior-superior aspect of the hip joint, and inserts on the greater trochanter of the femur above the insertion of the obturator internus muscle. Figure 5.30 and Table 5.1. A large part of the posterior lateral wall of the pelvic cavity is formed by the piriformis. In addition, this muscle separates the greater sciatic foramen into two regions, one above the muscle and one below. Vessels and nerves coursing between the pelvic cavity and the gluteal region pass through these two regions. Apertures in the pelvic wall. Each lateral pelvic wall has three major apertures through which structures pass between the pelvic cavity and other regions: the obturator canal, the greater sciatic foramen, and the lesser sciatic foramen. Obturator canal. At the top of the obturator foramen is the obturator canal, which is bordered by the obturator membrane, the associated obturator muscles, and the superior pubic ramus. Figure 5.3.1. The obturator nerve and vessels pass from the pelvic cavity to the thigh through this canal. Greater sciatic foramen. The greater sciatic foramen is a major route of communication between the pelvic cavity and the lower limb. Figure 5.1. It is formed by the greater sciatic notch in the pelvic bone, the sacrotuberous and the sacrospinous ligaments, and the spine of the ischium. The piriformis muscle passes through the greater sciatic foramen, dividing it into two parts. The superior gluteal nerves and vessels pass through the foramen above the piriformis. And passing through the foramen below the piriformis are the inferior gluteal nerves and vessels, the sciatic nerve, the pudendal nerve, the internal pudendal vessels, the posterior femoral cutaneous nerves, and the nerves to the obturator internus and quadratus femoris muscles. Lesser sciatic foramen. The lesser sciatic foramen is formed by the lesser sciatic notch of the pelvic bone, the ischial spine, the sacrospinous ligament, and the sacrotuberous ligament. Figure 5.3.1. The tendon of the obturator internus muscle passes through this foramen to enter the gluteal region of the lower limb. Figure 5.3.1. Apertures in the pelvic wall. Because the lesser sciatic foramen is positioned below the attachment of the pelvic floor, it acts as a route of communication between the perineum and the gluteal region. The pudendal nerve and internal pudendal vessels pass between the pelvic cavity above the pelvic floor and the perineum below the pelvic floor by first passing out of the pelvic cavity through the greater sciatic foramen and then looping around the ischial spine and sacrospinous ligament to pass through the lesser sciatic foramen to enter the perineum. The nerve to obturator internus follows a similar course. Pelvic outlet. The pelvic outlet is diamond-shaped, with the anterior part of the diamond defined predominantly by bone and the posterior part mainly by ligaments. Figure 5.32. In the midline anteriorly, the boundary of the pelvic outlet is the pubic symphysis. Extending laterally and posteriorly, the boundary on each side is the inferior border of the body of the pubis, the inferior ramus of the pubis, the ramus of the ischium, and the ischial tuberosity. Together, the elements on both sides form the pubic arch. From the ischial tuberosities, the boundaries continue posteriorly and medially along the sacrotuberous ligament on both sides to the coccyx. Terminal parts of the urinary and gastrointestinal tracts and the vagina pass through the pelvic outlet. The area enclosed by the boundaries of the pelvic outlet and below the pelvic floor is the perineum in the clinic. Pelvic measurements in obstetrics. Transverse and sagittal measurements of a woman's pelvic inlet and outlet can help in predicting the likelihood of a successful vaginal delivery. These measurements include the sagittal inlet between the promontory and the top of the pubic symphysis, the maximum transverse diameter of the inlet, the bispinous outlet, the distance between ischial spines and from the sagittal outlet, the distance between the tip of the coccyx and the inferior margin, the pubic symphysis. These measurements can be obtained using magnetic resonance imaging, which carries no radiation risk for the fetus or mother, figure 5.33. Pelvic floor. The pelvic floor is formed by the pelvic diaphragm and, in the anterior midline, the perineal membrane and the muscles in the deep perineal pouch. The pelvic diaphragm is formed by the levator ani and the coccygeus muscles from both sides. The pelvic floor separates the pelvic cavity above from the perineum below the pelvic diaphragm. The pelvic diaphragm is the muscular part of the pelvic floor, shaped like a bowl or funnel and attached superiorly to the pelvic walls. It consists of the levator ani and the coccygeus muscles, figure 5.34 and table 5.2. The pelvic diaphragm's circular line of attachment to the cylindrical pelvic wall passes on each side between the greater sciatic foramen and the lesser sciatic foramen. Thus, the greater sciatic foramen is situated above the level of the pelvic floor and is a route of communication between the pelvic cavity and the gluteal region of the lower limb, and Fig. 5.3. 3 sagittal T two-weighted magnetic resonance image of the lower abdomen and pelvis of a pregnant woman. The lesser sciatic foramen is situated below the pelvic floor, providing a route of communication between the gluteal region of the lower limb and the perineum. Levator ani. The 2 levator ani muscles originate from each side of the pelvic wall, course medially and inferiorly, and join together in the midline. The attachment to the pelvic wall follows the circular contour of the wall and includes the posterior aspect of the body of the pubic bone, a linear thickening called the tendinous arch in the fascia covering the obturator internus muscle, and the spine and ischium. At the midline, the muscles blend together posterior to the vagina in women and around the anal aperture in both sexes. Posterior to the anal aperture, the muscles come together as a ligament or rough called the anococcygeal ligament, anococcygeal body, and attaches to the coccyx. Anteriorly, the muscles are separated by a U-shaped. Table 5.2 muscles of the pelvic diaphragm, muscle levator ani coccygeus origin in a line around the pelvic wall beginning on the posterior aspect of the pubic bone and extending across the obturator internus muscle as a tendinous arch thickening of the obturator internus fascia to the ischial spine, and pelvic surface of the sacrospinous ligament insertion. The anterior part is attached to the superior surface of the perineal membrane. The posterior part meets its partner on the other side at the perineal body, around the anal canal, and along the anococcygeal ligament lateral margin of coccyx and related border of sacrum innervation branches, direct from the anterior ramus of S4, and by the inferior rectal branch of the pudendal nerves to the S4 branches from the anterior rami of S3 and S4 function contributes to the formation of the pelvic floor, which supports the pelvic viscera, maintains an angle between the rectum and anal canal, reinforces the external anal sphincter, and in women functions as a vaginal sphincter, contributes to the formation of the pelvic floor, which supports a defect or gap termed the urogenital hiatus. The margins of this hiatus merge with the walls of the associated viscera and with muscles in the deep perineal pouch below. The hiatus allows the urethra in both men and women, and the vagina in women, to pass through the pelvic diaphragm, Fig. 5.34. The levator ani muscles are divided into at least 3 collections of muscle fibers based on site of origin and relationship to viscera. In the midline, the pubococcygeus, the puborectalis, and the iliococcygeus muscles. The pubococcygeus originates from the body of the pubis and courses posteriorly to attach along the midline as far back as the coccyx. This part of the muscle is further subdivided on the basis of association with structures in the midline into the puboprostaticus, levator prostatae, the pubovaginalis, and the puboanalis muscles. A second major collection of muscle fibers, the puborectalis portion of the levator ani muscles, originates in association with the pubococcygeus muscle from the pubis and passes inferiorly on each side to form a sling around the terminal part of the gastrointestinal tract. This muscular sling maintains an angle or flexure, called a perineal flexure, at the anorectal junction. This angle functions as part of the mechanism that keeps the end of the gastrointestinal system closed. And the final part of the levator ani muscle is the iliococcygeus. This part of the muscle originates from the fascia that covers the obturator internus muscle. It joins the same muscle on the other side in the midline to form a ligament or raphe that extends from the anal aperture to the coccyx. The levator ani muscles help support the pelvic viscera and maintain closure of the rectum and vagina. They are innervated directly by branches from the anterior ramus of S4 and by branches of the pudendal nerves 2 to S4. Coccygeus. The two coccygeus muscles, one on each side, are triangular and overlie the sacrospinous ligaments. Together they complete the posterior part of the pelvic diaphragm, figure 5.4 and table 5.2. They are attached by their apices to the tips of the ischial spines and by their bases to the lateral margins of the coccyx and adjacent margins of the sacrum. The coccygeus muscles are innervated by branches from the anterior rami of S3 and S4 and participate in supporting the posterior aspect of the pelvic floor. In the clinic, defecation. At the beginning of defecation, closure of the larynx stabilizes the diaphragm and intra-abdominal pressure is increased by contraction of abdominal wall muscles. As defecation proceeds, the puborectalis muscle surrounding the anorectal junction relaxes, which straightens the anorectal angle. Both the internal and the external anal sphincters also relax to allow feces to move through the anal canal. Normally, the puborectal sling maintains an angle of about 90 degrees between the rectum and the anal canal and acts as a pinch valve to prevent defecation. When the puborectalis muscle relaxes, the anorectal angle increases to about 130 degrees to 140 degrees. The fatty tissue of the ischio-anal fossa allows for changes in the position and size of the anal canal and anus during defecation. During evacuation, the anorectal junction moves down and back, and the pelvic floor usually descends slightly. During defecation, the circular muscles of the rectal wall undergo a wave of contraction to push feces toward the anus. As feces emerge from the anus, the longitudinal muscles of the rectum and levator ani bring the anal canal back up. The feces are expelled, and the anus and rectum return to their normal positions. A magnetic resonance defecating proctogram is a fairly new imaging technique that allows assessment of different phases of defecation, including rectal function and behavior of the pelvic floor musculature during this process. It is useful in detecting pelvic organ abnormal descent, prolapse during dynamic scanning, and potential formation of cystocele or rectocele. Figure 5.35, Fig. 5.35 MRI defecating proctogram in sagittal plane showing active defecation. The perineal membrane and deep perineal pouch. The perineal membrane is a thick fascial triangular structure attached to the bony framework of the pubic arch. Figure 5.36a. It is oriented in the horizontal plane and has a free posterior margin. Anteriorly, there is a small gap, blue arrow in figure 5.36a, between the membrane and the inferior pubic ligament, a ligament associated with the pubic symphysis. The perineal membrane is related above to a thin space called the deep perineal pouch, deep perineal space Fig. 536b, which contains a layer of skeletal muscle and various neurovascular elements. The deep perineal pouch is open above and is not separated from more superior structures by a distinct layer of fascia. The part parts of the perineal membrane and structures in the deep perineal pouch, enclosed by the urogenital hiatus above, therefore contribute to the pelvic floor and support elements of the urogenital system in the pelvic cavity, even though the perineal membrane and deep perineal pouch are usually considered parts of the perineum. The perineal membrane and adjacent pubic arch provide attachment for the roots of the external genitalia, and the muscles associated with them. Figure 5.3.6c. The urethra penetrates vertically through a circular hiatus in the perineal membrane as it passes from the pelvic cavity above to the perineum below. In women, the vagina also passes through a hiatus in the perineal membrane just posterior to the urethral hiatus. Within the deep perineal pouch, a sheet of skeletal muscle functions as a sphincter, mainly for the urethra and as a stabilizer of the posterior edge of the perineal membrane. Figure 5.37 and Table 5.3. Anteriorly, a group of muscle fibers surround the urethra and collectively form the external urethral sphincter. And two additional groups of muscle fibers are associated with the urethra and vagina in women. One group forms the sphincter urethrovaginalis, which surrounds the urethra and vagina as a unit. The second group forms the compressor urethrae on each side, which originate from the ischiopubic rami and meet anterior to the urethra. Together with the external urethral sphincter, the sphincter urethrovaginalis and compressor urethrae facilitate closing of the urethra. In both men and women, a deep transverse perineal muscle on each side parallels the free margin of the perineal membrane and joins with its partner at the midline. These muscles are thought to stabilize the position of the perineal body, which is a midline structure along the posterior edge of the perineal membrane. Perineal body. The perineal body is an ill-defined but important connective tissue structure into which muscles of the pelvic floor and Figure 5.37 muscles in the deep perineal pouch, A in women, B in men. Table 5.3 muscles within the deep perineal pouch, muscle origin insertion, innervation function, external urethral from the inferior ramus, surrounds membranous part perineal branches of the compresses the membranous sphincter of the pubis on each side of urethra pudendal. Nerves 2 to S4 urethra relaxes during an adjacent walls of the micturition deep perineal pouch. Deep transverse medial aspect of ischioperineal body. Perineal branches of the stabilizes the position of the perineal ramus pudendal nerves 2 to S4 perineal body compressor urethrae ischiopubic ramus on blends with partner on other perineal branches of the functions as an accessory in women only, each side anterior to the urethra. Pudendal nerves 2 to S4 sphincter of the urethra sphincter perineal body passes forward lateral to the perineal branches of the functions as an accessory urethrovaginalis vagina to blend with partner pudendal nerves 2 to S4 sphincter of the urethra in women only on other side anterior to the also may facilitate closing urethra of the vagina. The perineum attach figure 5.38. It is positioned in the midline along the posterior border of the perineal membrane to which it attaches. The posterior end of the urogenital hiatus and the levator ani muscles is also connected to it. The deep transverse perineal muscles intersect at the perineal body. In women, the sphincter urethrovaginalis also attaches to the perineal body. Other muscles that connect to the perineal body include the external anal sphincter, the superficial transverse perineal muscles, and the bulbospongiosus muscles of the perineum. In the clinic, episiotomy. During childbirth, the perineal body may be stretched and torn. Traditionally, it was felt that if a perineal tear is likely, the obstetrician may proceed with an episiotomy. This is a procedure in which an incision is made in the perineal body to allow the head of the fetus to pass through the vagina. There are two types of episiotomies. A median episiotomy cuts through the perineal body, while a medial lateral episiotomy is an incision 45 degrees from the midline. The maternal benefits of this procedure have been thought to be less traumatic to the perineum and to result in decreased pelvic floor dysfunction after childbirth. However, more recent evidence suggests that an episiotomy should not be performed routinely. Review of data has failed to show a decrease in pelvic floor damage with routine use of episiotomies. Viscera. The pelvic viscera include parts of the gastrointestinal system, the urinary system, and the reproductive system. The viscera are arranged in the midline from front to back. The neurovascular supply is through branches that pass medially from vessels and nerves associated with the pelvic walls. Gastrointestinal system. Pelvic parts of the gastrointestinal system consist mainly of the rectum and the anal canal, although the terminal part of the sigmoid colon is also in the pelvic cavity, figure 539. Rectum. The rectum is continuous, above, with the sigmoid colon at about the level of vertebra C, and below with the anal canal as this structure penetrates the pelvic floor and passes through the perineum to end as the anus. The rectum, the most posterior element of the pelvic viscera, is immediately anterior to and follows the concave contour of the sacrum. The anorectal junction is pulled forward perineal flexure by the action of the puborectalis part of the levator ani muscle, so the anal canal moves in a posterior direction as it passes inferiorly through the pelvic floor. In addition to conforming to the general curvature of the sacrum in the anteroposterior plane, the rectum has three lateral curvatures, the upper and lower curvatures to the right and the middle curvature to the left. The lower part of the rectum is expanded to form the rectal ampulla. Finally, unlike the colon, the rectum lacks distinct taenia coli muscles, omental appendices, and saculations hostra of the colon, anal canal. The anal canal begins at the terminal end of the rectal ampulla, where it narrows at the pelvic floor. It terminates as the anus after passing through the perineum. As it passes through the pelvic floor, the anal canal is surrounded along its entire length by the internal and external anal sphincters, which normally keep it closed. The lining of the anal canal bears a number of characteristic structural features that reflect the proximate position of the anacoccygeal membrane in the fetus, which closes the terminal end of the developing gastrointestinal system in the fetus, and the transition from gastrointestinal mucosa to skin in the adult, figure 5.39b. The upper part of the anal canal is lined by mucosa similar to that lining the rectum, and is distinguished by a number of longitudinally oriented folds known as Fig. 5.39 rectum and anal canal. A. Left pelvic bone removed. B. Longitudinal section, anal columns, which are united inferiorly by crescentic folds termed anal valves. Superior to each valve is a depression termed an anal sinus. The anal valves together form a circle around the anal canal at a location known as the pectinate line, which marks the approximate position of the anal membrane in the fetus. Inferior to the pectinate line is a transition zone known as the anal pectin, which is lined by non-keratinized, stratified squamous epithelium. The anal pectin ends inferiorly at the anocutaneous line, white line, or where the lining of the anal canal becomes true skin. In the clinic, digital rectal examination. A digital rectal examination (DRE) is performed by placing the gloved and lubricated index finger into the rectum through the anus. The anal mucosa can be palpated for abnormal masses, and in women, the posterior wall of the vagina and the cervix can be palpated. In men, the prostate can be evaluated for any extraneous nodules or masses. In many instances, the digital rectal examination may be followed by proctoscopy or colonoscopy. An ultrasound probe may be placed into the rectum to assess the gynecological structures in females and the prostate in the male before performing a prostatic biopsy. A digital rectal examination also allows detection of fresh or altered blood in the rectum in patients with acute gastrointestinal bleeding or chronic anemia. Given the position of the colon and rectum in the abdominal pelvic cavity and its proximity to other organs, it is extremely important to accurately stage colorectal tumors. A tumor in the pelvis, for example, could invade the uterus or bladder. Assessing whether spread has occurred may involve ultrasound scanning, computed tomography, and magnetic resonance imaging. In the clinic, carcinoma of the colon and rectum. Carcinoma of the colon and rectum, colorectum, is a common and often lethal disease. Recent advances in surgery, radiotherapy, and chemotherapy have only slightly improved 5-year survival rates. The biological behavior of tumors of the colon and rectum is relatively predictable. Most of the tumors develop from benign polyps, some of which undergo malignant change. The overall prognosis is related to the degree of tumor penetration through the bowel wall and the presence or absence of lymphatic dissemination and the presence or absence of systemic metastases. Given the position of the colon and rectum in the abdominal pelvic cavity and its proximity to other organs, it is extremely important to accurately stage colorectal tumors. A tumor in the pelvis, for example, could invade the uterus or bladder. Assessing whether or not spread has occurred usually involves computed tomography assessment for distal metastases and magnetic resonance imaging local staging. Endoscopic ultrasound (EUS) is also used in some instances for local staging of rectal cancer. Urinary system. The pelvic parts of the urinary system consist of the terminal parts of the ureters, the bladder, and the proximal part of the urethra. Figure 5.40. Ureters. The ureters enter the pelvic cavity from the abdomen by passing through the pelvic inlet. On each side, the ureter crosses the pelvic inlet and enters the pelvic cavity in the area anterior to the bifurcation of the common iliac artery. From this point, it continues along the pelvic wall and floor to join the base of the bladder. In the pelvis, the ureter is crossed by ductus deferens in men and a uterine artery in women. In the clinic, iatrogenic injury of the ureters. Ureters can be injured during various surgeries within the abdomen and pelvis as they lie close to the dissection planes. The most common surgeries that can result in ureteric injury are total abdominal hysterectomy and bilateral salpingo-oophorectomy, removal of the uterus, fallopian tubes, and ovaries, laparoscopic vaginal hysterectomy, laparoscopic anterior resection of the rectum, and open left hemicolectomy. At increased risk of ureteric injury are patients with a bulky tumor, uterine, colonic, rectal, and those with a history of previous operations or pelvic irradiation, all of which make dissection of tissues more difficult. During surgery, the ureter can be crushed, cut open, devascularized, or avulsed. It can also be injured during cryoablation or electric cauterization to control intraoperative bleeding. Ureters can also undergo trauma during the course of ureteroscopy, a procedure where a small endoscope is introduced through the urethra and urinary bladder into one of the ureters to treat stones or tumors of the ureter, usually due to a tear or electrocauterization. Ureteric injury leads to high morbidity due to infection, and in most severe cases to renal impairment. The prognosis is improved when the diagnosis is made intraoperatively and the ureter is repaired immediately. Delayed diagnosis leads to urine leakage and contamination of the abdominal and pelvic cavity, development of sepsis, and in the case of injury near the vagina, a ureterovaginal fistula can develop. When the diagnosis is made postoperatively, sometimes diversion of urine flow is required and percutaneous nephrostomy is performed. Bladder. The bladder is the most interior element of the pelvic viscera. Although it is entirely situated in the pelvic cavity when empty, it expands superiorly into the abdominal cavity when full. Figure 5.40. The empty bladder is shaped like a three-sided pyramid that is tipped over to lie on one of its margins. Figure 5.41a. It has an apex, a base, superior surface, and two inferolateral surfaces. The apex of the bladder is directed toward the top of the pubic symphysis, a structure known as the median umbilical ligament A, Remnant of the embryological urachus that contributes to the formation of the bladder continues from it superiorly up the anterior abdominal wall to the umbilicus. The base of the bladder is shaped like an inverted triangle and faces posterior-inferiorly. The two ureters enter the bladder at each of the upper corners of the base, and the urethra drains inferiorly from the lower corner of the base. Inside, the mucosal lining on the base of the bladder is smooth and firmly attached to the underlying smooth muscle coat of the wall. Unlike elsewhere in the bladder where the mucosa is folded and loosely attached to the wall, the smooth, triangular area between the openings of the ureters and urethra on the inside of the bladder is known as the trigone, figure 5.41b. The inferolateral surfaces of the bladder are cradled between the levator ani muscles of the pelvic diaphragm and the adjacent obturator internus muscles above the attachment of the pelvic diaphragm. The superior surface is slightly domed. When the bladder is empty, it balloons upward as the bladder fills. Figure 5.41 bladder. A. Superolateral view. B. Trigone. Anterior view with the anterior part of the bladder cut away. Neck of bladder. The neck of the bladder surrounds the origin of the urethra at the point where the two inferolateral surfaces and the base intersect. The neck is the most inferior part of the bladder and also the most fixed part. It is anchored into position by a pair of tough fibromuscular bands which connect the neck and pelvic part of the urethra to the posterior-inferior aspect of each pubic bone. In women, these fibromuscular bands are termed pubovesical ligaments, figure 542a. Together with the perineal membrane and associated muscles, the levator ani muscles, and the pubic bones, these ligaments help support the bladder. In men, the paired fibromuscular bands are known as puboprostatic ligaments because they blend with the fibrous capsule of the prostate, which surrounds the neck of the bladder and adjacent part of the urethra, figure 542b. Although the bladder is considered to be pelvic in the adult, it has a higher position in children. At birth, the bladder is almost entirely abdominal. The urethra begins approximately at the upper margin of the pubic symphysis. With age, the bladder descends until after puberty when it assumes the adult position. Figure 5.42 ligaments that anchor the neck of the bladder and pelvic part of the urethra to the pelvic bones. A in women, B in men. In the clinic, bladder stones. In some patients, small calculi stones form in the kidneys. These may pass down the ureter, causing ureteric obstruction, and into the bladder, figure 543, where insoluble salts further precipitate on these small calculi to form larger calculi. Often these patients develop, or may already have, problems with bladder emptying, which leaves residual urine in the bladder. This urine may become infected, which alters the pH of the urine, permitting further precipitation of insoluble salts. If small enough, the stones may be removed via a transurethral route using specialized instruments. If the stones are too big, it may be necessary to make a suprapubic incision and enter the bladder retroperitoneally to remove them. Figure 5.43 intravenous urogram demonstrating a stone in the lower portion of the ureter. A. Control radiograph. B. Intravenous urogram post-micturition in the clinic. Suprapubic catheterization. In certain instances, it is necessary to catheterize the bladder through the anterior abdominal wall. For example, when the prostate is markedly enlarged and it is impossible to pass a urethral catheter, a suprapubic catheter may be placed. The bladder is a retroperitoneal structure and when full lies adjacent to the anterior abdominal wall. Ultrasound visualization of the bladder may be useful in assessing in the clinic, bladder cancer. Bladder cancer, figure 5.44, is the most common tumor of the urinary tract and is usually a disease of the 6th and 7th decades, although there is an increasing trend for younger patients to develop this disease. Approximately 1/3 of bladder tumors are multifocal. Fortunately, 2/3 are superficial tumors and amenable to local treatment. Bladder tumors may spread through the bladder wall and invade local structures, including the rectum, uterus in women, and lateral walls of the pelvic cavity. Prostatic involvement is not uncommon in male patients. The disease spreads via the internal iliac lymph nodes. Spread to distant metastatic sites rarely includes the lung. Large bladder tumors may produce complications, including invasion and obstruction of the ureters. Ureteric obstruction can then obstruct the kidneys and induce kidney failure. Moreover, bladder tumors can invade other structures of the pelvic cavity. Treatment for early-stage tumors includes local resection with preservation of the bladder. Diffuse tumors may be treated with local chemotherapy. More extensive tumors may require radical surgical removal of the bladder, cystectomy, and in men, the prostatectomy. Bladder reconstruction formation of so-called neobladder is performed in patients after cystectomy using part of a bowel, most commonly the ileum, urethra. The urethra begins at the base of the bladder and ends with an external opening in the perineum. The paths taken by the urethra differ significantly in women and men. In women, the urethra is short, being about 4 centimeters long. It travels a slightly curved course as it passes inferiorly through the pelvic floor into the perineum, where it passes. Size of this structure and, importantly, differentiating this structure from other potential abdominal masses. The procedure of suprapubic catheterization is straightforward and involves the passage of a small catheter on a needle in the midline, approximately 2 cm above the pubic symphysis. The catheter passes easily into the bladder without compromise of other structures and permits free drainage. Fig. 544 intravenous urogram, demonstrating a small tumor in the wall of the bladder through the deep perineal pouch and perineal membrane before opening in the vestibule that lies between the labia minora, figure 5.45a. The urethral opening is anterior to the vaginal opening in the vestibule. The inferior aspect of the urethra is bound at the anterior surface of the vagina. 2 small paraurethral mucus glands, Skene's glands, are associated with the lower end of the urethra. Each drains via a duct that opens onto the lateral margin of the external urethral orifice. Fig. In men, the urethra is long, about 20 centimeters, and bends twice along its course, figure 5.45b. Beginning at the base of the bladder and passing inferiorly through the prostate, it passes through the deep perineal pouch and perineal membrane and immediately enters the root of the penis. As the urethra exits the deep perineal pouch, it bends forward to course anteriorly in the root of the penis. When the penis is flaccid, the urethra makes another bend, this time inferiorly when passing from the root to the body of the penis. During erection, the bend between the root and body of the penis disappears. The urethra in men is divided into preprostatic, prostatic, membranous, and spongy parts. Preprostatic part. The preprostatic part of the urethra is about 1 centimeter long, extends from the base of the bladder to the prostate, and is associated with a circular cuff of smooth muscle fibers, the internal urethral sphincter. Contraction of this sphincter prevents retrograde movement of semen into the bladder during ejaculation. Prostatic part. The prostatic part of the urethra, figure 5.45c, is 3 to 4 centimeters long and is surrounded by the prostate. In this region, the lumen of the urethra is marked by a longitudinal midline fold of mucosa, the urethral crest. The depression on each side of the crest is the prostatic sinus. The ducts of the prostate empty into these 2 sinuses. Midway along its length, the urethral crest is enlarged to form a somewhat circular elevation, the seminal colliculus. In men, the seminal colliculus is used to determine the position of the prostate gland during transurethral transection of the prostate. A small blind-ended pouch, the prostatic utricle thought to be the homologue of the uterus in women, opens onto the center of the seminal colliculus. On each side of the prostatic utricle is the opening of the ejaculatory duct of the male reproductive system. Therefore, the connection between the urinary and reproductive tracts in men occurs in the prostatic part of the urethra, membranous part. The membranous part of the urethra is narrow and passes through the deep perineal pouch. Figure 5.45b. During its transit through this pouch, the urethra, in both men and women, is surrounded by skeletal muscle of the external urethral sphincter. Spongy urethra. The spongy urethra is surrounded by erectile tissue, the corpus spongiosum of the penis. It is enlarged to form a bulb at the base of the penis and again at the end of the penis to form the navicular fossa, figure 5.45b. The two bulbal urethral glands in the deep perineal pouch are part of the male reproductive system and open into the bulb of the spongy urethra. The external urethral orifice is the sagittal slit at the end of the penis. In the clinic, bladder infection. The relatively short length of the urethra in women makes them more susceptible than men to bladder infection. The primary symptom of urinary tract infection in women is usually inflammation of the bladder, cystitis. The infection can be controlled in most instances by oral antibiotics and, in the clinic, urethral catheterization. Urethral catheterization is often performed to drain urine from a patient's bladder when the patient is unable to micturate. When inserting urinary catheters, it is important to appreciate the gender anatomy of the patient. In men, the spongy urethra is surrounded by the erectile tissue of the bulb of the penis immediately inferior to the deep perineal pouch. The wall of this short segment of urethra is relatively thin and angles superiorly to pass through the deep perineal pouch. At this position, the urethra is vulnerable to damage, notably during cystoscopy. The membranous part of the urethra runs superiorly as it passes through the deep perineal pouch, resolves without complication. In children under 1 year of age, infection from the bladder may spread via the ureters to the kidneys, where it can produce renal damage and ultimately lead to renal failure. Early diagnosis and treatment are necessary. The prostatic part of the urethra takes a slight concave curve anteriorly as it passes through the prostate gland. In women, it is much simpler to pass catheters and cystoscopes because the urethra is short and straight. Urine may therefore be readily drained from a distended bladder without significant concern for urethral rupture. Occasionally, it is impossible to pass any form of instrumentation through the urethra to drain the bladder, usually because there is a urethral stricture or a prostatic enlargement. In such cases, an ultrasound of the lower abdomen will demonstrate a full bladder, figure 5.46, behind the anterior abdominal wall. A suprapubic catheter may be inserted into the bladder with minimal trauma through a small incision under local anesthetic. Reproductive system in men. The reproductive system in men has components in the abdomen, pelvis, and perineum. Figure 5.47a. The major components are testis, epididymis, ductus deferens, an ejaculatory duct on each side, and the urethra and penis in the midline. In addition, 3 types of accessory glands are associated with the system: on a single prostate, on a pair of seminal vesicles, and on a pair of bulbourethral glands. The design of the reproductive system in men is basically a series of ducts and tubules. The arrangement of parts and linkage to the urinary tract reflects its embryological development. Testes. The testes originally develop high on the posterior abdominal wall and then descend, normally before birth, through the inguinal canal in the anterior abdominal wall and into the scrotum of the perineum. During descent, the testes carry their vessels, lymphatics, and nerves, as well as their principal drainage ducts, the ductus deferens, vas deferens, with them. The lymph drainage of the testes is therefore to the lateral aortic or lumbar nodes and preaortic nodes in the abdomen, and not to the inguinal or pelvic lymph nodes. Each ellipsoid-shaped testis is enclosed within the end of an elongated musculofascial pouch, which is continuous with the anterior abdominal wall and projects into the scrotum. The spermatic cord is the tube-shaped connection between the pouch in the scrotum and the abdominal wall. The sides and anterior aspect of the testis are covered by a closed sac of peritoneum, the tunica vaginalis, which originally connected to the abdominal cavity. Normally after testicular descent, the connection closes, leaving a fibrous remnant. Each testis, figure 5.47b, is composed of seminiferous tubules and interstitial tissue surrounded by a thick connective tissue capsule, the tunica albuginea. Spermatozoa are produced by the seminiferous tubules. The 400 to 600 highly coiled seminiferous tubules are modified at each end to become straight tubules which connect to a collecting chamber. The rete testis is in a thick, vertically oriented linear wedge of connective tissue, the mediastinum testis, projecting from the capsule into the posterior aspect of the gonad. Approximately 12 to 20 efferent ductules originate from the upper end of the rete testis, penetrate the capsule, and connect with the epididymis. In the clinic, testicular tumors. Tumors of the testis account for a small percentage of malignancies in men. However, they generally occur in younger patients between 20 and 40 years of age. When diagnosed at an early stage, most of these tumors are curable by surgery and chemotherapy. Early diagnosis of testicular tumors is extremely important. Abnormal lumps can be detected by palpation, and diagnosis can be made using ultrasound. Simple ultrasound scanning can reveal the extent of the local tumor, usually at an early stage. Surgical removal of the malignant testis is often carried out using an inguinal approach. The testis is not usually removed through a scrotal incision because it is possible to spread tumor cells into the subcutaneous tissues of the scrotum, which has a different lymphatic drainage than the testis. In the clinic, ectopic testes. Interrupted descent of testis leads to an empty scrotal sac and abnormal location of the testis, which can lie anywhere along the usual route of descent. Most commonly, the testis is present in the inguinal canal, where it can be palpated. This condition is usually diagnosed at birth or within the first year of life. A higher incidence of ectopic undescended testis occurs in premature births, 30% than in term births, 3-5, and normally the ectopic testis can complete its descent within the first 3 months after a child is born. Therefore, watchful waiting is recommended for the first couple of months. A specialist referral is usually made at 6 months if the testis is still absent from the scrotal sac. It is crucial to make the diagnosis early so that an appropriate management plan can be initiated to avoid or reduce the risk of complications such as testicular malignancy, subfertility or infertility, testicular torsion, and inguinal hernia due to patent processus vaginalis. If surgical correction is required, the ectopic testis is moved from the inguinal canal into the scrotum orchiopexy. During mobilization of the testis, dissection of tissues must be performed carefully to avoid injuring the ilioinguinal nerve adjacent to the spermatic cord. At the time of orchiopexy, the patent processus vaginalis is closed and any inguinal hernia, if present, is repaired. Epididymis. The epididymis courses along the posterolateral side of the testis, figure 5.47b. It has 2 distinct components, and the efferent ductules, which form an enlarged coiled mass that sits on the posterior superior pole of the testis and forms the head of the epididymis, and the true epididymis, which is a single, long coiled duct into which the efferent ductules all drain and which continues inferiorly along the posterolateral margin of the testis as the body of the epididymis and enlarges to form the tail of the epididymis at the inferior pole of the testis. During passage through the epididymis, spermatozoa acquire the ability to move and fertilize an egg. The epididymis also stores spermatozoa until ejaculation. The end of the epididymis is continuous with the ductus deferens. Ductus deferens. The ductus deferens is a long muscular duct that transports spermatozoa from the tail of the epididymis in the scrotum to the ejaculatory duct in the pelvic cavity, figure 5.47a. It ascends in the scrotum as a component of the spermatic cord and passes through the inguinal canal in the anterior abdominal wall. After passing through the deep inguinal ring, the ductus deferens bends medially around the lateral side of the inferior epigastric artery and crosses the external iliac artery and the external iliac vein at the pelvic inlet to enter the pelvic cavity. The duct descends medially on the pelvic wall, deep to the peritoneum, and crosses the ureter posterior to the bladder. It continues inframedially along the base of the bladder, anterior to the rectum, almost to the midline, where it is joined by the duct of the seminal vesicle to form the ejaculatory duct. Between the ureter and ejaculatory duct, the ductus deferens expands to form the ampulla of the ductus deferens. The ejaculatory duct penetrates through the prostate gland to connect with the prostatic urethra. In the clinic, vasectomy. The ductus deferens transports spermatozoa from the tail of the epididymis in the scrotum to the ejaculatory duct in the pelvic cavity. Because it has a thick, smooth muscle wall, it can be easily palpated in the spermatic cord between the testes and the superficial inguinal ring. Also, because it can be accessed through skin and superficial fascia, it is amenable to surgical dissection and surgical division. When this is carried out bilaterally, vasectomy, patient is rendered sterile. This is a useful method for male contraception. Seminal vesicle. Each seminal vesicle is an accessory gland of the male reproductive system that develops as a blind-ended tubular outgrowth from the ductus deferens, figure 5.47a. The tube is coiled with numerous pocket-like outgrowths and is encapsulated by connective tissue to form an elongate, structure situated between the bladder and rectum. The seminal vesicle is immediately lateral to and follows the course of the ductus deferens at the base of the bladder. The duct of the seminal vesicle joins the ductus deferens to form the ejaculatory duct, figure 5.48. Secretions from the seminal vesicle contribute significantly to the volume of the ejaculate semen, prostate. The prostate is an unpaired accessory structure of the male reproductive system that surrounds the urethra and the pelvic cavity, figs 5.47a and 5.48. It lies immediately inferior to the bladder, posterior to the pubic symphysis, and anterior to the rectum. The prostate is shaped like an inverted rounded cone with a larger base, which is continuous above with the neck of the bladder, and a narrower apex, which rests below on the pelvic floor. The inferolateral surfaces of the prostate are in contact with the levator ani muscles that together cradle the prostate between them. The prostate develops as 30 to 40 individual complex glands, which grow from the urethral epithelium into the surrounding wall of the urethra. Collectively, these glands enlarge the wall of the urethra into what is known as the prostate. However, the individual glands retain their own ducts, which empty independently into the prostatic sinuses on the posterior aspect of the urethral lumen. See figure 5.45c. Secretions from the prostate, together with secretions from the seminal vesicles, contribute to the formation of semen during ejaculation. The ejaculatory ducts pass almost vertically in an antero-inferior direction through the posterior aspect of the prostate to open into the prostatic urethra. Bulbourethral glands. The bulbourethral glands, see figure 5.47a, one on each side, are small pea-shaped mucus glands situated within the deep perineal pouch. They are lateral to the membranous part of the urethra. The duct from each gland passes inframedially through the perineal membrane to open into the bulb of the spongy urethra at the root of the penis. Together with small glands positioned along the length of the spongy urethra, the bulbourethral glands contribute to lubrication of the urethra and the pre-ejaculatory emission from the penis. In the clinic, prostate problems. Prostate cancer is one of the most commonly diagnosed malignancies in men, and often the disease is advanced at diagnosis. Prostate cancer typically occurs in the peripheral zone of the prostate, see figure 5.48, and is relatively asymptomatic. In many cases, it is diagnosed by a digital rectal examination, DRE, figure 5.49a, and by blood tests, which include serum acid phosphatase and serum prostate-specific antigen PSA. In rectal exams, the tumor's prostate feels rock hard. The diagnosis is usually made by obtaining a number of biopsies of the prostate. Ultrasound is used during the biopsy procedure to image the prostate for the purpose of taking measurements and for needle placement. Ultrasound can also be used to aid planning radiotherapy by placing special metal markers called fiducials under direct ultrasound guidance through the rectal wall into or near the tumor. This allows maximization of the radiation dose to the tumor while protecting healthy tissue. Benign prostatic hypertrophy is a disease of the prostate that occurs with increasing age in most men, figure 5.49b. It generally involves the more central regions of the prostate, see figure 5.48, which gradually enlarge. The prostate feels bulky on Dre. Owing to the more central hypertrophic change of the prostate, the urethra is compressed and a urinary outflow obstruction develops in a number of patients. With time, the bladder may become hypertrophied in response to the urinary outflow obstruction. In some male patients, the obstruction becomes so severe that urine cannot be passed and transurethral or suprapubic catheterization is necessary. Despite being a benign disease, benign prostatic hypertrophy can therefore have a marked effect on the daily lives of many patients. Figure 5.49 axial T, two-weighted magnetic resonance images of prostate problems. A small prostatic cancer in the peripheral zone of a normal-sized prostate. B, benign prostatic hypertrophy in women. The reproductive tract in women is contained mainly in the pelvic cavity and perineum, although during pregnancy the uterus expands into the abdominal cavity. Major components of the system consist of an ovary on each side, a uterus, vagina, and clitoris in the midline, figure 5.50. In addition, a pair of accessory glands, the greater vestibular glands, are associated with the tract. Ovaries. Like the testes in men, the ovaries develop high on the posterior abdominal wall and then descend before birth, bringing with them their vessels, lymphatics, and nerves. Unlike the testes, the ovaries do not migrate through the inguinal canal into the perineum, but stop short and assume a position on the lateral wall of the pelvic cavity, figure 5.51. The ovaries are the sites of egg production, oogenesis. Mature eggs are ovulated into the peritoneal cavity and normally directed into the adjacent openings of the uterine tubes by cilia on the ends of the uterine tubes. The ovaries lie adjacent to the lateral pelvic wall, just inferior to the pelvic inlet. Each of the two almond-shaped ovaries is about 3 centimeters long and is suspended by a mesentery, the mesovarium, that is a posterior extension of the broad ligament, figure 5.51 ovaries, and broad ligament. In the clinic, ovarian cancer. Ovarian cancer remains one of the major challenges in oncology. The ovaries contain numerous cell types, all of which can undergo malignant change and require different imaging and treatment protocols, and ultimately have different prognoses. Ovarian tumors most commonly originate from the ovarian surface germinal epithelium that is continuous at a sharp transition zone with the peritoneum of the mesovarium. Many factors have been linked with the development of ovarian tumors, including a strong family history. Ovarian cancer may occur at any age, but more typically it occurs in older women. Cancer of the ovaries may spread via the blood and lymphatics, and frequently metastasizes directly into the peritoneal cavity. Such direct peritoneal cavity spread allows the passage of tumor cells along the paracolic gutters and over the liver, from where this disease may disseminate easily. Unfortunately, many patients already have metastatic and diffuse disease, figure 5.52 at the time of diagnosis. In the clinic, imaging the ovaries can be visualized using ultrasound. If the patient drinks enough water, the bladder becomes enlarged and full. This fluid-filled cavity provides an excellent acoustic window, behind which the uterus and ovaries may be identified by transabdominal scanning with ultrasound. This technique also allows obstetricians and technicians to view a fetus and record its growth throughout pregnancy. Some patients are not suitable for transabdominal scanning, in which case a probe may be passed into the vagina, permitting close visualization of the uterus, the contents of the rectouterine pouch of Douglas, and the ovaries. The ovaries can also be visualized laparoscopically. Many countries have introduced screening programs for cervical cancer where women are regularly called for smear tests. Uterus. The uterus is a thick-walled muscular organ in the midline between the bladder and rectum. See figure 5.51. It consists of a body and a cervix, and inferiorly, it joins the vagina, figure 5.53. Superiorly, uterine tubes project laterally from the uterus and open into the peritoneal cavity immediately adjacent to the ovaries. Figure 5.52, sagittal magnetic resonance image demonstrating ovarian cancer. Figure 5.53, uterus, anterior view. The anterior halves of the uterus and vagina have been cut away. The body of the uterus is flattened anteroposteriorly and above the level of origin of the uterine tubes. Figure 5.53 has a rounded superior end fundus of the uterus. The cavity of the body of the uterus is a narrow slit when viewed laterally and is shaped like an inverted triangle when viewed anteriorly. Each of the superior corners of the cavity is continuous with the lumen of a uterine tube. The inferior corner is continuous with the central canal of the cervix. Implantation of the blastocyst normally occurs in the body of the uterus. During pregnancy, the uterus dramatically expands superiorly into the abdominal cavity. In the clinic, hysterectomy. A hysterectomy is the surgical removal of the uterus. This is usually complete excision of the body, fundus, and cervix of the uterus, though occasionally the cervix may be left in situ. In some instances, the uterine fallopian tubes and ovaries are removed as well. This procedure is called a total abdominal hysterectomy and bilateral salpingo-oophorectomy. Hysterectomy, oophorectomy, and salpingo-oophorectomy may be performed in patients who have reproductive malignancy, such as uterine, cervical, and ovarian cancers. Other indications include a strong family history of reproductive disorders, endometriosis, and excessive bleeding. Occasionally, the uterus may need to be removed postpartum because of excessive postpartum bleeding. A hysterectomy is performed through a transverse suprapubic incision, Pfannenstiel's incision. During the procedure, tremendous care is taken to identify the distal ureters and to ligate the nearby uterine arteries without damage to the ureters. Uterine tubes. The uterine tubes extend from each side of the superior end of the body of the uterus to the lateral pelvic wall and are enclosed within the upper margins of the mesosalpinx portions of the broad ligaments CP 477. Because the ovaries are suspended from the posterior aspect of the broad ligaments, the uterine tubes pass superiorly over and terminate laterally to the ovaries. Each uterine tube has an expanded trumpet-shaped end, the infundibulum, which curves around the superlateral pole of the related ovary, figure 5.54. The margin of the infundibulum is rimmed with small finger-like projections termed fimbria. The lumen of the uterine tube opens into the peritoneal cavity at the narrowed end of the infundibulum. Medial to the infundibulum, the tube expands to form the ampulla and then narrows to form the isthmus before joining with the body of the uterus. The fimbriated infundibulum facilitates the collection of ovulated eggs from the ovary. Fertilization normally occurs in the ampulla. In the clinic, tubal ligation. After ovulation, the unfertilized egg is gathered by the fimbriae of the uterine tube. The egg passes into the uterine tube, where it is normally fertilized in the ampulla. The zygote then begins development and passes into the uterine cavity, where it implants in the uterine wall. A simple and effective method of birth control is to surgically clip the uterine tubes, preventing spermatozoa from reaching the ovum. This simple short procedure is performed under general anesthetic. A small laparoscope is passed into the peritoneal cavity, and special equipment is used to identify the tubes. Cervix. The cervix forms the inferior part of the uterus and is shaped like a short, broad cylinder with a narrow central channel. The body of the uterus normally arches forward anti-flexed on the cervix over the superior surface of the emptied bladder, figure 5.55a. In addition, the cervix is angled forward, anteverted on the vagina, so that the inferior end of the cervix projects into the upper anterior aspect of the vagina. Because the end of the cervix is dome-shaped, it bulges into the vagina, and a gutter, or fornix, is formed around the margin of the cervix where it joins the vaginal wall, figure 5.55b. The tubular central canal of the cervix opens, below as the external OS, into the vaginal cavity, and above as the internal OS, into the uterine cavity, fig. 555 uterus and vagina. A. Angles of anteflexion and anteversion. B. The cervix protrudes into the vagina. In the clinic, carcinoma of the cervix and uterus. Carcinoma of the cervix, figure 5.56, and uterus is a common disease. Diagnosis is by inspection, cytology, examination of the cervical cells, imaging, biopsy, and dilation and curettage danza of the uterus. Carcinoma of the cervix and uterus may be treated by local resection, removal of the uterus, hysterectomy, and adjuvant chemotherapy. The tumor spreads via lymphatics to the internal and common iliac lymph nodes. Many countries have introduced screening programs for cervical cancer where women are regularly called for smear tests. The age of women included in the screening population varies depending on the country. Figure 5.56, picture taken through a speculum inserted into the vagina demonstrating cervical cancer. See figure 5.84E on P. 519 for a view of the normal cervix. Vagina. The vagina is the copulatory organ in women. It is a distensible fibromuscular tube that extends from the perineum through the pelvic floor and into the pelvic cavity. Figure 5.57 vagina. A. Left half of pelvis cut away. B. Vaginal fornices and cervix as viewed through a speculum. Figure 5.57a. The internal end of the canal is enlarged to form a region called the vaginal vault. The anterior wall of the vagina is related to the base of the bladder and to the urethra. In fact, the urethra is embedded in or fused to the anterior vaginal wall. Posteriorly, the vagina is related principally to the rectum. Inferiorly, the vagina opens into the vestibule of the perineum immediately posterior to the external opening of the urethra. From its external opening, the introitus, the vagina courses posterior-superiorly through the perineal membrane and into the pelvic cavity where it is attached by its anterior wall to the circular margin of the cervix. The vaginal fornix is the recess formed between the margin of the cervix and the vaginal wall. Based on position, the fornix is subdivided into a posterior fornix, an anterior fornix, and two lateral fornices, fig. 557a and C fig. 555. The vaginal canal is normally collapsed so that the anterior wall is in contact with the posterior wall. By using a speculum to open the vaginal canal, a physician can see the domed inferior end of the cervix, the vaginal fornices, and the external OS of the cervical canal in a patient figure 5.57b. During intercourse, semen is deposited in the vaginal vault. Spermatozoa make their way into the external OS of the cervical canal, pass through the cervical canal into the uterine cavity, and then continue through the uterine cavity into the uterine tubes where fertilization normally occurs in the ampulla, or fascia. Fascia in the pelvic cavity lines the pelvic walls, surrounds the bases of the pelvic viscera, and forms sheaths around blood vessels and nerves that course medially from the pelvic walls to reach the viscera in the midline. This pelvic fascia is a continuation of the extraperitoneal connective tissue layer found in the abdomen. In women, a rectovaginal septum separates the posterior surface of the vagina from the rectum, figure 5.58a. Condensations of fascia form ligaments that extend from the cervix to the anterior pubocervical ligament, lateral transverse cervical or cardinal ligament, and posterior uterosacral ligament pelvic walls, 558a. These ligaments, together with the perineal membrane, the levator ani muscles, and the perineal body are thought to stabilize the uterus in the pelvic cavity. The most important of these ligaments are the transverse cervical or cardinal ligaments, which extend laterally from each side of the cervix and vaginal vault to the related pelvic wall in the clinic. The recto-uterine pouch. The recto-uterine pouch of Douglas, is an extremely important clinical region situated between the rectum and uterus. When the patient is in the supine position, the recto-uterine pouch is the lowest portion of the abdominopelvic cavity and is a site where infection and fluids typically collect. It is impossible to palpate this region transabdominally, but it can be examined by transvaginal and transrectal digital palpation. If an abscess is suspected, it may be drained through the vagina or the rectum without necessitating transabdominal surgery. In men, a condensation of fascia around the anterior and lateral region of the prostate, prostatic fascia, contains and surrounds the prostatic plexus of veins and is continuous posteriorly with the rectovesical septum, which separates the posterior surface of the prostate and base of the bladder from the rectum. Figure 5.58b. Peritoneum. The peritoneum of the pelvis is continuous at the pelvic inlet with the peritoneum of the abdomen. In the pelvis, the peritoneum drapes over the pelvic viscera in the midline, forming and pouches between adjacent viscera and folds and ligaments between viscera and pelvic walls. Anteriorly, median and medial umbilical folds of peritoneum cover the embryological remnants of the urachus and umbilical arteries, respectively. Figure 5. These folds ascend out of the pelvis and onto the anterior abdominal wall. Posteriorly, peritoneum drapes over the anterior and lateral aspects of the upper third of the rectum, but only the anterior surface of the middle third of the rectum is covered by peritoneum. The lower third of the rectum is not covered at all in women. In women, the uterus lies between the bladder and rectum, and the uterine tubes extend from the superior aspect of the uterus to the lateral pelvic walls, figure 559a. As a consequence, a shallow vesicouterine pouch occurs anteriorly between the bladder and uterus, and a deep rectouterine pouch of Douglas's occurs posteriorly between the uterus and rectum. In addition, a large fold of peritoneum, the broad ligament, with a uterine tube enclosed in its superior margin and an ovary attached posteriorly, is located on each side of the uterus and extends to the lateral pelvic walls. In the midline, the peritoneum descends over the posterior surface of the uterus and cervix and onto the vaginal wall adjacent to the posterior vaginal fornix. It then reflects onto the anterior and lateral walls of the rectum. The deep pouch of peritoneum formed between the anterior surface of the rectum and posterior surfaces of the uterus, cervix, and vagina is the rectouterine pouch. A sharp sickle-shaped ridge of peritoneum recturine fold occurs on each side near the base of the rectouterine pouch. The rectouterine folds overlie the uterosacral ligaments, which are condensations of pelvic fascia that extend from the cervix to the posterolateral pelvic walls. Broad ligament. The broad ligament is a sheet-like fold of peritoneum, oriented in the coronal plane that runs from the lateral pelvic wall to the uterus, and encloses a uterine tube in its superior margin and suspends the ovary from its posterior aspect, figure 5.59a. The uterine arteries cross the ureters at the base of the broad ligaments, and the ligament of the ovary and round ligament of the uterus are enclosed within the parts of the broad ligament related to ovary and uterus, respectively. The broad ligament has three parts: mesometrium, the largest part of the broad ligament, which extends from the lateral pelvic walls to the body of the uterus; then the mesosalpinx, the most superior part of the broad ligament, which suspends the uterine tube in the pelvic cavity; and the mesovarium, a posterior extension of the broad ligament, which attaches to the ovary. The peritoneum of the mesovarium is continuous with the ovarian surface germinal epithelium, see figure 5.59a insert. The ovaries are positioned with their long axis in the vertical plane. The ovarian vessels, nerves, and lymphatics enter the superior pole of the ovary from a lateral position and are covered by another raised fold of peritoneum, which with the structures it contains forms the suspensory ligament of the ovary infundibulopelvic ligament. The inferior pole of the ovary is attached to a fibromuscular band of tissue, the ligament of the ovary, which courses medially in the margin of the mesovarium to the uterus, and then continues anterolaterally as the round ligament of the uterus, figure 5.59a. The round ligament of the uterus passes over the pelvic inlet to reach the deep inguinal ring, and then courses through the inguinal canal to end in connective tissue related to the labium majus in the perineum. Both the ligament of the ovary and the round ligament of the uterus are remnants of the gubernaculum, which attaches the gonad to the labioscrotal swellings in the embryo in men. In men, the visceral peritoneum drapes over the top of the bladder onto the superior poles of the seminal vesicles, and then reflects onto the anterior and lateral surfaces of the rectum, figure 5.59b. A rectovesical pouch occurs between the bladder and rectum. Nerves, somatic plexuses, sacral and coccygeal plexuses. The sacral and coccygeal plexuses are situated on the posterolateral wall of the pelvic cavity and generally occur in the plane between the muscles and blood vessels. They are formed by the ventral rami of S1 to Keo, with a significant contribution from L4 and L5, which enter the pelvis from the lumbar plexus, figure 5.60. Nerves from these mainly somatic plexuses contribute to the innervation of the lower limb and muscles of the pelvis and perineum. Cutaneous branches supply skin over the medial side of the foot, the posterior aspect of the lower limb, and most of the perineum. Figure 5.60 sacral and coccygeal plexuses. Sacral plexus. The sacral plexus on each side is formed by the anterior rami of S1 to S4 and the lumbosacral trunk L4 and L5, figure 5. The plexus is formed in relation to the anterior surface of the piriformis muscle, which is part of the posterolateral pelvic wall. Sacral contributions to the plexus pass out of the anterior sacral foramina and course laterally and inferiorly on the pelvic wall. The lumbosacral trunk, consisting of part of the anterior ramus of L4 and all of the anterior ramus of L5, courses vertically into the pelvic cavity from the abdomen by passing immediately anterior to the sacroiliac joint. Gray rami communicantes from ganglia of the sympathetic trunk connect with each of the anterior rami and carry postganglionic sympathetic fibers destined for the figure 5.6. One components and branches of the sacral and coccygeal plexuses. Periphery to the somatic nerves, figure 5.62. In addition, special visceral nerves, pelvic splanchnic nerves, originating from S2 to S4, deliver preganglionic parasympathetic fibers to the pelvic part of the prevertebral plexus figs, 5.60 and 5.61. Each anterior ramus has ventral and dorsal divisions that combine with similar divisions from other levels to form terminal nerves, figure. The anterior ramus of S4 has only a ventral division. Branches of the sacral plexus include the sciatic nerve and gluteal nerves, which are major nerves of the lower limb, and the pudendal nerve, which is the nerve of the perineum, table 5.4. Numerous smaller branches supply the pelvic wall, floor, and lower limb. Most nerves originating from the sacral plexus leave the pelvic cavity by passing through the greater sciatic foramen, inferior to the piriformis muscle, and enter the gluteal region of the lower limb. Other nerves leave the pelvic cavity using different routes. A few nerves do not leave the pelvic cavity and course directly into the muscles in the pelvic cavity. Finally, two nerves that leave the pelvic cavity through the greater sciatic foramen loop around the ischial spine and sacrospinous ligament, and pass medially through the lesser sciatic foramen to supply structures in the perineum and lateral pelvic wall. Sciatic nerve. The sciatic nerve is the largest nerve of the body and carries contributions from L4 to S3 figs 5.60 and 5.61. It unforms on the anterior surface of the piriformis muscle and leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis. Two sympathetic trunks in the punks in the pelvis. Sacral plexus, sciatic spinal segments, L4 to S3 motor function, all muscles in the posterior or hamstring compartment of the thigh, including the hamstring part of the adductor magnuses. Except for the short head of the biceps, all muscles in the posterior compartment of the leg. All muscles in the sole of the foot, sensory cutaneous function. Skin on posterolateral and lateral surfaces of foot and sole of foot. Tibial part L4 to S2 motor function, short head of biceps in the posterior compartment of the thigh, all muscles in the anterior, and lateral compartments of the leg extensor digitorum brevis in the foot, also contributes to the supply of the first dorsal interosseous muscle, sensory cutaneous function skin on the anterolateral surface of the leg and dorsal surface of the foot. Common fibular part S2 to S4 motor function, skeletal muscles in the perineum, including the external urethral and anal sphincters and levator ani, overlaps in supply of the levator ani and external sphincter with branches directly from ventral division of S4 sensory cutaneous function, most skin of the perineum, penis and clitoris, pudendal L4 to S1 motor function, gluteus medius, gluteus minimus and tensor fasciae latae superior gluteal L5 to S2 motor function, gluteus maximus inferior gluteal L5 to S2 motor function, obturator internus and superior gemellus nerve to obturator internus and superior gemellus. Table 5.4. Branches of the sacral and coccygeal plexuses. Spinal segments in parentheses do not consistently participate. Contate branch L4 to S1 motor function, quadratus femoris and inferior gemellus. Nerve to quadratus femoris and inferior gemellus S1. S3 sensory cutaneous function skin on the posterior aspect of the thigh, posterior femoral cutaneous, posterior cutaneous nerve of thigh S2. S3 sensory cutaneous function skin over gluteal fold, overlaps with posterior femoral cutaneous, perforating cutaneous S1, S2, motor function piriformis muscle nerve to piriformis nerves to levator ani, coccygeus and external anal sphincter pelvic splanchnic nerves, coccygeal plexus S4, S2, S3, 4, S4 to co-motor function levator ani, coccygeus and external anal sphincter, overlaps with pudendal nerve. Sensory cutaneous function, small patch of skin between anus and coccyx, motor, visceral function. Visceral motor, preganglionic, parasympathetic to pelvic part of prevertebral plexus, stimulate erection, modulate mobility in, gastrointestinal system, distal to the left colic flexure, inhibitory to internal urethral sphincter, sensory visceral function, visceral afferents that follow the parasympathetics from pelvic viscera and distal parts of colon. Pain from cervix, and possibly from bladder and proximal urethra, sensory cutaneous function, perianal skin, passes through the gluteal region into the thigh, where it divides into its two major branches, the common fibular nerve, common peroneal nerve, and the tibial nerve. Dorsal divisions of L4, L5, S1, and S2 are carried in the common fibular part of the nerve, and the ventral divisions of L4, L5, S1, S2, and S3 are carried in the tibial part. Innervates muscles in the posterior compartment of the thigh, and muscles in the leg and foot, and carries sensory fibers from the skin of the foot and lateral leg. Pudendal nerve. The pudendal nerve forms anteriorly to the lower part of the piriformis muscle from ventral divisions of S2 to S4 figs, 5.6 or figs 6.1. It leaves the pelvic cavity through the greater sciatic foramen, inferior to the piriformis muscle, and enters the gluteal region and courses into the perineum by immediately passing around the sacrospinous ligament, where the ligament joins the ischial spine, and through the lesser sciatic foramen. This course takes the nerve out of the pelvic cavity around the peripheral attachment of the pelvic floor and into the perineum, and is accompanied throughout its course by the internal pudendal vessels and innervates the skin and skeletal muscles of the perineum, including the external anal and external urethral sphincters. In the clinic, pudendal block. Pudendal block anesthesia is performed to relieve the pain associated with childbirth. Although the use of this procedure is less common since the widespread adoption of epidural anesthesia, it provides an excellent option for women who have a contraindication to neuraxial anesthesia, e.g., spinal anatomy, low platelets, too close to delivery. Pudendal blocks are also used for certain types of chronic pelvic pain and in some rectal or urological procedures. The injection is usually given where the pudendal nerve crosses the lateral aspect of the sacrospinous ligament near its attachment to the ischial spine. During childbirth, a finger inserted into the vagina can palpate the ischial spine. The needle is passed transcutaneously to the medial aspect of the ischial spine and around the sacrospinous ligament. Infiltration is performed and the perineum is anesthetized. Pudendal nerve blocks can also be performed with imaging guidance using fluoroscopy, computed tomography, or ultrasound to localize the nerve rather than relying purely on anatomical landmarks. Other branches of the sacroplexus. Other branches of the sacroplexus include in motor branches to muscles of the gluteal region, pelvic wall, and pelvic floor, superior and inferior gluteal nerves, nerve 2, obturator internus and superior gemellus, nerve to quadratus femoris and inferior gemellus, nerve to piriformis, nerves to levator ani, and sensory nerves to skin over the inferior gluteal region and posterior aspects of the thigh and upper leg, perforating cutaneous nerve and posterior cutaneous nerve of the thigh, FIGS 5.6 high, FIG 6.1. The superior gluteal nerve, formed by branches from the dorsal divisions of L4 to S1, leaves the pelvic cavity through the greater sciatic foramen superior to the piriformis muscle and supplies muscles in the gluteal region, gluteus medius, gluteus minimus, and tensor fasciae latae, tensor fasciae lata muscles. The inferior gluteal nerve, formed by branches from the dorsal divisions of L5 to S2, leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle and supplies the gluteus maximus, the largest muscle in the gluteal region. Both superior and inferior gluteal nerves are accompanied by corresponding arteries. The nerve to the obturator internus and the associated superior gemellus muscle originates from the ventral divisions of L5 to S2 and leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle. Like the pudendal nerve, it passes around the ischial spine and through the lesser sciatic foramen to enter the perineum and supply the obturator internus muscle from the medial side of the muscle, inferior to the attachment of the levator ani muscle, the nerve to the quadratus femoris muscle, and the inferior gemellus muscle, and the posterior cutaneous nerve of the thigh, posterior femoral cutaneous nerve also. Leave the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle and course to muscles and skin respectively in the lower limb. Unlike most of the other nerves originating from the sacral plexus, which leave the pelvic cavity through the greater sciatic foramen either above or below the piriformis muscle, the perforating cutaneous nerve leaves the pelvic cavity by penetrating directly through the sacrotuberous ligament and then courses to skin over the inferior aspect of the buttocks. The nerve to the piriformis and a number of small nerves to the levator ani and coccygeus muscles originate from the sacral plexus and pass directly into their target muscles without leaving the pelvic cavity. The obturator nerve L2 to L4 is a branch of the lumbar plexus. It passes inferiorly along the posterior abdominal wall within the psoas muscle, emerges from the medial surface of the psoas, passes posteriorly to the common iliac artery and medially to the internal iliac artery at the pelvic inlet, and then courses along the lateral pelvic wall. It leaves the pelvic cavity by traveling through the obturator canal and supplies the adductor region of the thigh. Coccygeal plexus. The small coccygeal plexus has a minor contribution from S4 and is formed mainly by the anterior rami of S5 and CO, which originate inferiorly to the pelvic floor. They penetrate the coccygeus muscle to enter the pelvic cavity and join with the anterior ramus of S4 to form a single trunk from which small anacoccygeal nerves originate, table 5.4. These nerves penetrate the muscle in the overlying sacrospinous and sacrotuberous ligaments and pass superficially to innervate skin in the anal triangle of the perineum. Visceral plexuses. Paravertebral sympathetic chain. The paravertebral part of the visceral nervous system is represented in the pelvis by the inferior ends of the sympathetic trunks, figure 5.63a. Each trunk enters the pelvic cavity from the abdomen by passing over the ALA of the 486 figure 5.63 pelvic extensions of the prevertebral plexus. A. Anterior view. Figure 5.63, Con B. Enter medial view of right side of plexus. Sacrum medially to the lumbosacral trunks and posteriorly to the iliac vessels. The trunks course inferiorly along the anterior surface of the sacrum, where they are positioned medially to the anterior sacral foramina. 4 ganglia occur along each trunk, anteriorly to the coccyx, the 2. Trunks join to form a single small terminal ganglion, the ganglion impar. The principal function of the sympathetic trunks in the pelvis is to deliver postganglionic sympathetic fibers to the anterior rami of sacral nerves for distribution to the periphery, mainly to parts of the lower limb and perineum. This is accomplished by gray rami communicantes, which connect the trunks to the sacral anterior rami. In addition to gray rami communicantes, other branches, the sacral splanchnic nerves, join and contribute to the pelvic part of the prevertebral plexus associated with innervating pelvic viscera, figure 5.63a, pelvic extensions of the prevertebral plexus. The pelvic parts of the prevertebral plexus carry sympathetic, parasympathetic, and visceral afferent fibers, figure 5.63a. Pelvic parts of the plexus are associated with innervating pelvic viscera and erectile tissues of the perineum. The prevertebral plexus enters the pelvis as 2 hypogastric nerves, one on each side, that cross the pelvic inlet medially to the internal iliac vessels, figure 5.63a. The hypogastric nerves are formed by the separation of the fibers in the superior hypogastric plexus into right and left bundles. The superior hypogastric plexus is situated anterior to vertebra LV between the promontory of the sacrum and the bifurcation of the aorta. When the hypogastric nerves are joined by pelvic splanchnic nerves carrying preganglionic parasympathetic fibers from S2 to S4, the pelvic plexuses, inferior hypogastric plexuses, are formed, figure 5.63. The inferior hypogastric plexuses, one on each side, course in an inferior direction around the pelvic walls, medially to major vessels and somatic nerves. They give origin to the following subsidiary plexuses, which innervate the pelvic viscera: the rectal plexus, the uterovaginal plexus, the prostatic plexus, and the vesical plexus. Terminal branches of the inferior hypogastric plexuses penetrate and pass through the deep perineal pouch and innervate erectile tissues of the penis and the clitoris in the perineum, figure 5.63b. In men, these nerves, called cavernous nerves, are extensions of the prostatic plexus. The pattern of distribution of similar nerves in women is not entirely clear, but they are likely extensions of the uterovaginal plexus. Sympathetic fibers. Sympathetic fibers enter the inferior hypogastric plexuses from the hypogastric nerves and from branches, sacral splanchnic nerves, of the upper sacral parts of the sympathetic trunks, figure 5.63a. Ultimately, These nerves are derived from preganglionic fibers that leave the spinal cord in the anterior roots, mainly of T10 to L2. These fibers innervate blood vessels, and cause contraction of smooth muscle in the internal urethral sphincter in men and the internal anal sphincters in both men and women, can cause smooth muscle contraction associated with the reproductive tract and with the accessory glands of the reproductive system, and are important in moving secretions from the epididymis and associated glands into the urethra to form semen during ejaculation. Parasympathetic fibers. Parasympathetic fibers enter the pelvic plexus and pelvic splanchnic nerves that originate from spinal cord levels S2 to S4, figure 5.6, 3a. They are generally vasodilatory, stimulate bladder contraction, stimulate erection, and modulate activity of the enteric nervous system of the colon distal to the left colic flexure. In addition to pelvic viscera, some of the fibers from the pelvic plexus course superiorly in the prevertebral plexus or as separate nerves and pass into the inferior mesenteric plexus of the abdomen. Visceral afferent fibers. Visceral afferent fibers follow the course of the sympathetic and parasympathetic fibers to the spinal cord. Afferent fibers that enter the cord in lower thoracic levels and lumbar levels with sympathetic fibers generally carry pain. However, pain fibers from the cervix and some pain fibers from the bladder and urethra may accompany parasympathetic nerves to sacral levels of the spinal cord. In the clinic, prostatectomy and impotence. It may be necessary to perform radical surgery to cure cancer of the prostate. To do this, the prostate and its attachments around the base of the bladder, including the seminal vesicles, must be removed en masse. Parts of the inferior hypogastric plexus in this region give rise to nerves that innervate the erectile tissues of the penis. Impotence may occur if these nerves cannot be or are not preserved during removal of the prostate. For the same reasons, women may experience sexual dysfunction if similar nerves are damaged during pelvic surgery, for example, during a total hysterectomy. In the clinic, robotic prostatectomy. This is a new and innovative way of performing radical prostatectomy in patients with prostate cancer. The patient is placed on an operating table near a so-called patient unit consisting of a high-resolution camera and 3 arms containing microsurgical instruments. The surgeon operates the robot from a computer console and views the surgical field on a monitor as magnified 3D images. The operator, blood vessels, arteries. The major artery of the pelvis and perineum is the internal iliac artery on each side, figure 5.64. In addition to providing a blood supply to most of the pelvic viscera, pelvic usually makes a number of incisions between 1 centimeter to 2 centimeters wide, through which the camera and surgical instruments are inserted into the pelvis. The surgeon's hand movements are filtered and translated by the robot into very fine and precise movements of the micro tools. This markedly increases the precision of prostate removal and reduces the risk of nerve damage and potential development of post-surgical erectile dysfunction. Walls and floor and structures in the perineum, including erectile tissues of the clitoris and the penis. This artery gives rise to branches that follow nerves into the gluteal region of the lower limb. Other vessels that originate in the abdomen and contribute to the supply of pelvic structures include the median sacral artery and, in women, the ovarian arteries. Internal iliac artery. The internal iliac artery originates from the common iliac artery on each side, approximately at the level of the intervertebral disc between LV and SI, and lies anteromedial to the sacroiliac joint, figure 5.64. The vessel courses inferiorly over the pelvic inlet, and then divides into anterior-posterior trunks at the level of the superior border of the greater sciatic foramen. Branches from the posterior trunk contribute to the supply of the lower posterior abdominal wall, the posterior pelvic wall, and the gluteal region. Branches from the interior trunk supply the pelvic viscera, the perineum, the gluteal region, the adductor region of the thigh, and in the fetus, the placenta. Posterior trunk Branches of the posterior trunk of the internal iliac artery are the iliolumbar artery, the lateral sacral artery, and the superior gluteal artery, figure 5.64. The iliolumbar artery ascends laterally back out of the pelvic inlet and divides into a lumbar branch and an iliac branch. The lumbar branch contributes to the supply of the posterior abdominal wall, psoas and quadratus lumborum muscles, and coda equina via a small spinal branch that passes through the intervertebral foramen between LV and C. The iliac branch passes laterally into the iliac fossa to supply muscle and bone. The lateral sacral arteries, usually two, originate from the posterior division of the internal iliac artery and course medially and inferiorly along the posterior pelvic wall. They give rise to branches that pass into the anterior sacral foramina to supply related bone and soft tissues, structures in the vertebral, sacral canal, and skin and muscle posterior to the sacrum. The superior gluteal artery is the largest branch of the internal iliac artery and is the terminal continuation of the posterior trunk. It courses posteriorly, usually passing between the lumbosacral trunk and anterior ramus of S1, to leave the pelvic cavity through the greater sciatic foramen above the piriformis muscle and enter the gluteal region of the lower limb. This vessel makes a substantial contribution to the blood supply of muscles and skin in the gluteal region, and also supplies branches to adjacent muscles and bones of the pelvic walls. Anterior trunk. Branches of the anterior trunk of the internal iliac artery include the superior vesical artery, the umbilical artery, the inferior vesical artery, the middle rectal artery, the uterine artery, the vaginal artery, the obturator artery, the internal pudendal artery, and the inferior gluteal artery, figure 5.65. The first branch of the anterior trunk is the umbilical artery, which gives origin to the superior vesical artery and then travels forward just inferior to the margin of the pelvic inlet. Anteriorly, the vessel leaves the pelvic cavity and ascends on the internal aspect of the anterior abdominal wall to reach the umbilicus. In the fetus, the umbilical artery is large and carries blood from the fetus to the placenta. After birth, the vessel closes distally to the origin of the superior vesical artery and eventually becomes a solid fibrous cord. On the anterior abdominal wall, the cord raises a fold of peritoneum termed the medial umbilical fold. The fibrous remnant of the umbilical artery itself is the medial umbilical ligament. The superior vesical artery normally originates from the root of the umbilical artery and courses medially and inferiorly to supply the superior aspect of the bladder and distal parts of the ureter. In men, it also may give rise to an artery that supplies the ductus deferens. In the inferior vesical artery occurs in men and supplies branches to the bladder, ureter, seminal vesicle, and prostate. The vaginal artery in women is the equivalent of the inferior vesical artery in men, and descending to the vagina, supplies branches to the vagina and to adjacent parts of the bladder and rectum. The vaginal artery and uterine artery may originate together as a common branch from the anterior trunk, or the vaginal artery may arise independently. The middle rectal artery courses medially to supply the rectum. The vessel anastomoses with the superior rectal artery, which originates from the inferior mesenteric artery in the abdomen, and the inferior rectal artery, which originates from the internal pudendal artery in the perineum. The obturator artery courses anteriorly along the pelvic wall and leaves the pelvic cavity via the obturator canal, together with the obturator nerve above and figure 5.6. 5 branches of the anterior trunk of the internal iliac artery. A male. Obturator vein below it enters and supplies the adductor region of the thigh. The internal pudendal artery courses inferiorly from its origin in the anterior trunk and leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle. In association with the pudendal nerve on its medial side, the vessel passes laterally to the ischial spine and then through the lesser sciatic foramen to enter the perineum. The internal pudendal artery is the main artery of the perineum. among the structures it supplies are the erectile tissues of the clitoris and the penis. The inferior gluteal artery is a large terminal branch of the anterior trunk of the internal iliac artery. It passes between the anterior rami S1 and S2 or S2 and S3 of the sacral plexus and leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle. It enters and contributes to the blood supply of the gluteal region and anastomoses with a network of vessels around the hip joint. A uterine artery in women courses medially and anteriorly in the base of the broad ligament to reach the cervix figs, 5.65 billions and 5.66. Along its course, the vessel crosses the ureter and passes superiorly to the lateral vaginal fornix. Once the vessel reaches the cervix, it ascends along the lateral margin of the uterus to reach the uterine tube, where it curves laterally and anastomoses with the ovarian artery. The uterine artery is the major blood supply to the uterus and enlarges significantly during pregnancy. Through anastomosis with other arteries, the vessel contributes to the blood supply of the ovary and vagina as well, ovarian arteries. In women, the gonadal ovarian vessels originate from the abdominal aorta and then descend across the pelvic inlet and supply the ovaries. Anastomose with terminal parts of the uterine arteries, Fig. 5.66. On each side, the vessels travel in the suspensory ligament of the ovary, the infundibulopelvic ligament, as they cross the pelvic inlet to the ovary. Branches pass through the mesovarium to reach the ovary and through the mesometrium of the broad ligament to anastomose with the uterine artery. The ovarian arteries enlarge significantly during pregnancy to augment the uterine blood supply. Median sacral artery. The median sacral artery, Figs. 5.6, 5a, and 5.66, originates from the posterior surface of the aorta, just superior to the aortic bifurcation at vertebral level in the abdomen. It descends in the midline, crosses the pelvic inlet, and then courses along the anterior surface of the sacrum and coccyx. It gives rise to the last pair of lumbar arteries and to branches that anastomose with the iliolumbar and lateral sacral arteries. Figure 5.66 uterine and vaginal arteries. Veins. Pelvic veins follow the course of all branches of the internal iliac artery except for the umbilical artery and the iliolumbar artery, figure 5.67a. On each side, the veins drain into internal iliac veins, which leave the pelvic cavity to join common iliac veins situated just superior and lateral to the pelvic inlet. Within the pelvic cavity, extensive interconnected venous plexuses are associated with the surfaces of the viscera, bladder, rectum, prostate, uterus, and vagina. Together, these plexuses form the pelvic plexus of veins. The part of the venous plexus surrounding the rectum and anal canal drains via superior rectal veins, tributaries of inferior mesenteric veins into the hepatic portal system, and via middle and inferior rectal veins into the caval system. This pelvic plexus is an important porticable shunt when the hepatic portal system is blocked. Figure 5.67b. The inferior part of the rectal plexus around the anal canal has two parts, an internal and an external. The internal rectal plexus is in connective tissue between the internal anal sphincter and the epithelium lining the canal. This plexus connects superiorly with longitudinally arranged branches of the superior rectal vein that lie 1. Figure 5.67 pelvic veins, A, in a man with the left side of the pelvis and most of the viscera removed. B, veins associated with the rectum and anal canal in each anal column. When enlarged, these branches form varices or internal hemorrhoids, which originate above the pectinate line and are covered by colonic mucosa. The external rectal plexus circles the external anal sphincter and is subcutaneous. Enlargement of vessels in the external rectal plexus results in external hemorrhoids. The single deep dorsal vein that drains erectile tissues of the clitoris and the penis does not follow branches of the internal pudendal artery into the pelvic cavity. Instead, this vein passes directly into the pelvic cavity through a gap formed between the arcuate pubic ligament and the anterior margin of the perineal membrane. The vein joins the prostatic plexus of veins in men and the vesical bladder plexus of veins in women. Superficial veins that drain the skin of the penis and corresponding regions of the clitoris drain into the external pudendal veins, which are tributaries of the great saphenous vein in the thigh. In addition to tributaries of the internal iliac vein, median sacral veins and ovarian veins parallel the courses of the median sacral artery and ovarian artery, respectively, and leave the pelvic cavity to join veins in the abdomen. The median sacral veins coalesce to form a single vein that joins either the left common iliac vein or the junction of the two common iliac veins to form the inferior vena cava. The ovarian veins follow the course of the corresponding arteries. On the left, they join the left renal vein, and on the right, they join the inferior vena cava in the abdomen. Lymphatics. Lymphatics from most pelvic viscera drain mainly into lymph nodes distributed along the internal iliac and external iliac arteries, and their associated branches Fig 568, which drain into nodes associated with the common iliac arteries, and then into the lateral aortic or lumbar nodes associated with the lateral surfaces of the abdominal aorta. In turn, these lateral aortic or lumbar nodes drain into the lumbar trunks, which continue to the origin of the thoracic duct at approximately vertebral level TXII. Lymphatics from the ovaries and related parts of the uterus and uterine tubes leave the pelvic cavity superiorly and drain via vessels that accompany the ovarian arteries directly into lateral aortic or lumbar nodes and, in some cases, into the pre-aortic nodes on the anterior surface of the aorta. In addition to draining pelvic viscera, nodes along the internal iliac artery also receive drainage from the gluteal region of the lower limb and from deep areas of the perineum. The perineum is a diamond-shaped region positioned inferiorly to the pelvic floor between the thighs. Its peripheral boundary is the pelvic outlet. Its ceiling is the pelvic diaphragm, the levator ani, and coccygeus muscles, and its narrow lateral. Walls are formed by the walls of the pelvic cavity below the attachment of the levator ani muscle, figure 5.69a. The perineum is divided into an interior urogenital triangle and a posterior anal triangle. The urogenital triangle is associated with the openings of the urinary systems and the reproductive systems and functions to anchor the external genitalia. The anal triangle contains the anus and the external anal sphincter. The pudendal nerve S2 to S4 and the internal pudendal artery are the major nerve and artery of the region. Borders and ceiling. The margin of the perineum is marked by the inferior border of the pubic symphysis at its anterior point, the tip of the coccyx at its posterior point, and the ischial tuberosities at each of the lateral points, figure 5.69a. The lateral margins are formed by the ischiopubic rami anteriorly and by the sacrotuberous ligaments posteriorly. The pubic symphysis, the ischial tuberosities, and the coccyx can be palpated on the patient. The perineum is divided into two triangles by an imaginary line between the two ischial tuberosities and figure 5.69a. Anterior to the line is the urogenital triangle, and posterior to the line is the anal triangle. Significantly, the two triangles are not in the same plane. In the anatomical position, the urogenital triangle is oriented in the horizontal plane, whereas the anal triangle is tilted upward at the transtubercular line so that it faces more posteriorly. The roof of the perineum is formed mainly by the levator ani muscles that separate the pelvic cavity above from the perineum below. These muscles, one on each side, form a cone or funnel-shaped pelvic diaphragm with the anal aperture at its inferior apex in the anal triangle. Anteriorly, in the urogenital triangle, a U-shaped defect in the muscles, the urogenital hiatus, allows the passage of the urethra and vagina. Perineal membrane and deep perineal pouch. The perineal membrane CPP 449 to 451, is a thick fiber sheet that fills the urogenital triangle, figure 5.69b. It has a free posterior border, which is anchored in the midline to the perineal body and is attached laterally to the pubic arch. Immediately superior to the perineal membrane is a thin region termed the deep perineal pouch, containing a layer of skeletal muscle and neurovascular tissues. Among the skeletal muscles in the pouch, CP 451, figure 537, is the external urethral sphincter. The perineal membrane and deep perineal pouch provide support for the external genitalia, which are attached to its inferior surface. Also, the parts of the perineal membrane and deep perineal pouch inferior to the urogenital hiatus in the levator ani provide support for the pelvic viscera above the urethra, leaves the pelvic cavity, and enters the perineum by passing through the deep perineal pouch and perineal membrane. In women, the vagina also passes through these structures posterior to the urethra, ischio-anal fossae and their anterior recesses. Because the levator ani muscles course medially from their origin on the lateral pelvic walls above to the anal aperture and urogenital hiatus below, inverted wedge-shaped gutters occur between the levator ani muscles and adjacent pelvic walls as the two structures diverge inferiorly, figure 5.70. In the anal triangle, these gutters, one on each side of the anal aperture, are termed ischio-anal fossae. The lateral wall of each fossa is formed mainly by the ischium, obturator internus muscle, and sacrotuberous ligament. The medial wall is the levator ani muscle. The medial and lateral walls converge superiorly where the levator ani muscle attaches to the fascia overlying the obturator internus muscle. The ischio-anal fossae allow movement of the pelvic diaphragm and expansion of the anal canal during defecation. The ischio-anal fossae of the anal triangle are continuous anteriorly with recesses that project into the urogenital triangle superior to the deep perineal pouch. These anterior recesses of the ischio-anal fossae are shaped like three-sided pyramids that have been tipped onto one of their sides, figure 5.70c. The apex of each pyramid is closed and points anteriorly toward the pubis. The base is open and continuous posteriorly with its related ischio-anal fossa. The inferior wall of each pyramid is the deep perineal pouch. The superomedial wall is the levator ani muscle, and the superolateral wall is formed mainly by the obturator internus muscle. The ischio-anal fossae and their anterior recesses are normally filled with fat. In the clinic, abscesses in the ischio-anal fossae. The anal mucosa is particularly vulnerable to injury and may be easily torn by hard feces. Occasionally, patients develop inflammation and infection of the anal canal sinuses or crypts. This infection can spread between the sphincters, producing intersphincteric fistulas. The infection can track superiorly into the pelvic cavity or laterally into the ischio-anal fossae. Anal triangle. The anal triangle of the perineum faces posterior-inferiorly and is defined laterally by the medial margins of the sacrotuberous ligaments, anteriorly by a horizontal line between the two ischial tuberosities, and posteriorly by the coccyx. The ceiling of the anal triangle is the pelvic diaphragm, which is formed by the levator ani and coccygeus muscles. The anal aperture occurs centrally in the anal triangle and is related on either side to an ischio-anal fossa. The anal triangle of the perineum faces posterior-inferiorly and is defined laterally by the medial margins of the sacrotuberous ligaments, anteriorly by a horizontal line between the two ischial tuberosities, and posteriorly by the coccyx. The ceiling of the anal triangle is the pelvic diaphragm, which is formed by the levator ani and coccygeus muscles. The anal aperture occurs centrally in the anal triangle and is related on either side to an ischio-anal fossa. The major muscle in the anal triangle is the external anal sphincter. The external anal sphincter, which surrounds the anal canal, is formed by skeletal muscle and consists of three parts: deep, superficial, and subcutaneous. Arranged sequentially along the canal from superior to inferior, figure 5.69b, table 5.5. The deep part is a thick ring-shaped muscle that circles the upper part of the anal canal and blends with the fibers of the levator ani muscle. The superficial part also surrounds the anal canal, but is anchored anteriorly to the perineal body and posteriorly to the coccyx and anococcygeal ligament. The subcutaneous part is a horizontally flattened disc of muscle that surrounds the anal aperture just beneath the skin. The external anal sphincter is innervated by inferior rectal branches of the pudendal nerve and by branches directly from the anterior ramus of S4. In the clinic, hemorrhoids. A hemorrhoid is an engorgement of the venous plexus at or inside the anal sphincter. It is a common complaint and has prevalence of approximately 4% in the United States. Hemorrhoids have a slight genetic predisposition, however. Straining during bowel movements, obesity, and sedentary lifestyle can also produce hemorrhoids. The symptoms include irritation, pain, and swelling. Hemorrhoids occurring at the anal verge, distal boundary of the anal canal, are typically called external hemorrhoids. Internal hemorrhoids occur inside the rectum and have a tendency to bleed. Prolapsed hemorrhoids are internal hemorrhoids that pass outside the anal canal and form lumps, which may undergo thrombosis and become painful. There are many treatments for hemorrhoids, which include ligation above the pectinate dentate line using simple rubber bands or surgical excision. Surgery to this region is not without complications, and care must be taken to preserve the internal anal sphincter. In the back of every physician's mind is the concern that the rectal bleeding or symptoms may not be attributable to hemorrhoids. Therefore, excluding a tumor within the bowel is as important as treating the hemorrhoids. Urogenital triangle. The urogenital triangle of the perineum is the anterior half of the perineum and is oriented in the horizontal plane. It contains the roots of the external genitalia, figure 5.71, and the openings of the urogenital system. The urogenital triangle is defined laterally by the ischiopubic rami and posteriorly by an imaginary line between the ischial tuberosities and anteriorly by the inferior margin of the pubic symphysis. As with the anal triangle, the roof or ceiling of the urogenital triangle is the levator ani muscle. Unlike the anal triangle, the urogenital triangle contains a strong fibromuscular support platform. The perineal membrane and deep perineal pouch, CPP 449 to 451, which is attached to the pubic arch. Anterior extensions of the ischio-anal fossae occur between the deep perineal pouch and the levator ani muscle on each side. Between the perineal membrane and the membranous layer of superficial fascia is the superficial perineal pouch. The principal structures in this pouch are the erectile tissues of the penis and clitoris and associated skeletal muscles. Structures in the superficial perineal pouch. The superficial perineal pouch contains erectile structures that join together to form the penis in men and the clitoris in women, and skeletal muscles that are associated mainly with parts of the erectile structures attached to the perineal membrane and adjacent bone. Each erectile structure consists of a central core of expandable vascular tissue and its surrounding connective tissue capsule. Erectile tissues. Two sets of erectile structures join to form the penis and the clitoris. A pair of cylindrically shaped corpora cavernosa, one on each side of the urogenital triangle, are anchored by their proximal ends to the pubic arch. These attached parts are often termed the crura, from the Latin for legs of the clitoris or the penis. The distal ends of the corpora, which are not attached to bone, form the body of the clitoris in women and the dorsal parts of the body of the penis in men. The second set of erectile tissue surrounds the openings of the urogenital system. In women, a pair of erectile structures termed the bulbs of the vestibule are situated, one on each side, at the vaginal opening and are firmly anchored to the perineal membrane, Fig. 571a. Small bands of erectile tissues connect the anterior ends of these bulbs to a single small P-shaped erectile mass, the glans, clitoris, which is positioned in the midline at the end of the body of the clitoris and anterior to the opening of the urethra. In men, a single large erectile mass, the corpus spongiosum, is the structural equivalent to the bulbs of the vestibule, the glans clitoris, and the interconnecting bands of erectile tissues in women, figure 5.71b. The corpus spongiosum is anchored at its base to the perineal membrane. Its proximal end, which is not attached, forms the ventral part of the body of the penis and expands over the end of the body of the penis to form the glans penis. This pattern in men results from the absence of a vaginal opening and from the fusion of structures across the midline during embryological development. As the originally paired erectile structures fuse, they enclose the urethral opening and form an additional channel that ultimately becomes most of the penile part of the urethra. As a consequence of this fusion and growth in men, the urethra is enclosed by the corpus spongiosum and opens at the end of the symphyg penis. This is unlike the situation in women, where the urethra is not enclosed by erectile tissue of the clitoris and opens directly into the vestibule of the perineum, clitoris. The clitoris is composed of two corpora cavernosa and the glans clitoris, figure 5.71a. As in the penis, it has an attached part root and a free part body. Unlike the root of the penis, the root of the clitoris technically consists only of the two crura. Although the bulbs of the vestibule are attached to the glans clitoris by thin bands of erectile tissue, they are not included in the attached part of the clitoris. The body of the clitoris, which is formed only by the unattached parts of the two corpora cavernosa, angles posteriorly and is embedded in the connective tissues of the perineum. The body of the clitoris is supported by a suspensory ligament that attaches superiorly to the pubic symphysis. The glans clitoris is attached to the distal end of the body and is connected to the bulbs of the vestibule by small bands of erectile tissue. The glans clitoris is exposed in the perineum, and the body of the clitoris can be palpated through skin. Penis. The penis is composed mainly of the two corpora cavernosa and the single corpus spongiosum, which contains the urethra, figure 5.71b. As in the clitoris, it has an attached part root and a free part body. And the root of the penis consists of the two crura, which are proximal parts of the corpora cavernosa attached to the pubic arch, and the bulb of the penis, which is the proximal part of the corpus spongiosum, anchored to the perineal membrane. The body of the penis, which is covered entirely by skin, is formed by the tethering of the two proximal free parts of the corpora cavernosa and the related free part of the corpus spongiosum. The base of the body of the penis is supported by two ligaments, the suspensory ligament of the penis attached superiorly to the pubic symphysis, and the more superficially positioned fundiform ligament of the penis attached above to the linea alba of the anterior abdominal wall and split below into two bands that pass on each side of the penis and unite inferiorly. Because the anatomical position of the penis is erect, the paired corpora are defined as dorsal in the body of the penis and the single corpus spongiosum as ventral, even though the positions are reversed in the non-erect flaccid penis. The corpus spongiosum expands to form the head of the penis glans penis over the distal ends of the corpora cavernosa fig. 571b. Erection. Erection of the penis and clitoris is a vascular event generated by parasympathetic fibers carried in pelvic splanchnic nerves from the anterior rami of S2 to S4, which enter the inferior hypogastric part of the prevertebral plexus and ultimately pass through the deep perineal pouch and perineal membrane to innervate the erectile tissues. Stimulation of these nerves causes specific arteries in the erectile tissues to relax. This allows blood to fill the tissues, causing the penis and clitoris to become erect. Arteries supplying the penis and clitoris are branches of the internal pudendal artery. Branches of the pudendal. Nerves 2 to S4 carry general sensory nerves from the penis and clitoris. Greater vestibular glands. The greater vestibular glands, Bartholin's glands, are seen in women. They are small pea-shaped mucus glands that lie posterior to the bulbs of the vestibule on each side of the vaginal opening, and are the female homologs of the bulbourethral glands in men, figure 5.7. However, the bulbourethral glands are located within the deep perineal pouch, whereas the greater vestibular glands are in the superficial perineal pouch. The duct of each greater vestibular gland opens into the vestibule of the perineum along the posterolateral margin of the vaginal opening. Like the bulbourethral glands in men, the greater vestibular glands produce secretion during sexual arousal. Muscles. The superficial perineal pouch contains 3 pairs of muscles, the ischiocavernosus, bulbospongiosus, and superficial transverse perineal muscles, figure 5.72 and table 5.6. 2 of these 3 pairs of muscles are associated with the roots of the penis and clitoris. The other pair is associated with the perineal body. Ischiocavernosus. The 2 ischiocavernosus muscles cover the crura of the penis and clitoris, fig 572. Each muscle is anchored to the medial margin of the ischial tuberosity and related ischial ramus, and passes forward to attach to the sides and inferior surface of the related crus, and forces blood from the crus into the body of the erect penis and clitoris. Bulbospongiosus. The 2 bulbospongiosus muscles are associated mainly with the bulbs of the vestibule in women, and with the attached part of the corpus spongiosum in men, figure 5. In women, each bulbospongiosus muscle is anchored posteriorly to the perineal body and courses anterolaterally over the inferior surface of the related greater vestibular gland and the bulb of the vestibule to attach to the surface of the bulb and to the perineal membrane, fig 572a. Other fibers course anterolaterally to blend with the fibers of the ischiocavernosus muscle, and still others travel anteriorly and arch over the body of the clitoris. In men, the bulbospongiosus muscles are joined in the midline to a raphe on the inferior surface of the bulb of the penis. The raphe is anchored posteriorly to the perineal body. Muscle fibers course anterolaterally on each side from the raphe and perineal body to cover each side of the suspensory ligament of clitoris. Table 5.6. Muscles of the superficial perineal pouch. Muscles origin, insertion, innervation function. Ischiocavernosus. Ischiotuberosity, crus of penis and clitoris pudendal nerve move blood from crura into the and ramus 2 to S4 body of the erect penis and clitoris. Bulbospongiosus in women, perineal body in women. Bulbovestibule, pudendal nerve move blood from attached parts of in men. Perineal body, perineal membrane, body of S2 to S4, the clitoris and penis into the glands midline raphe clitoris, and corpus cavernosum in men, removal of residual urine in men, bulbospongiosis from urethra after urination, perineal membrane, corpus pulsatile emission of semen during cavernosum ejaculation, superficial ischiotuberosity, perineal body, pudendal nerve stabilize the perineal body transverse and removes 2 to S4 perineal. Bulb of the penis and attached to the perineal membrane and connective tissue of the bulb. Others extend anterolaterally to associate with the crura and attach anteriorly to the ischiocavernosus muscles. In both men and women, the bulbospongiosus muscles compress attached parts of the erect corpus spongiosum and bulbs of the vestibule and force blood into more distal. In the clinic, emission and ejaculation of semen. In men, emission is the formation of semen, and ejaculation is the expulsion of semen from the penis. Although erection of the penis is a vascular event generated by parasympathetic nerves from spinal levels S to S4, the formation of semen in the urethra is caused by the contraction of smooth muscle of the ducts and glands of the reproductive system that is innervated by the sympathetic part of the visceral nervous system. Ejaculation of semen from the penis is through the action of skeletal muscles innervated by somatic motor nerves, smooth muscle in the duct system of the male reproductive tract and in the accessory glands is innervated by sympathetic fibers from the lower thoracic and upper lumbar spinal levels, T12, L1, 2. The fibers pass in the clinic. Erectile dysfunction. Erectile dysfunction, ED, is a complex condition in which men are unable to initiate or maintain penile erection. When this affects erections during sleep and with self-stimulation as well as with a partner, vascular and/or nerve impairment is present. This generalized type of ED increases with age and is recognized as a risk factor for coronary artery disease. It is frequently associated with cardiovascular disease, diabetes, and neurological conditions including Parkinson's disease, spinal cord injuries, multiple sclerosis, and as nerve damage from pelvic surgeries or radiation for pelvic malignancies. Low testosterone states can impair erections and consistently prevent sleep-induced erections. Medications including serotonin reuptake inhibitors, SSRIs, thiazides, and anti-androgens can also underlie ED. When only partnered erections are problematic, psychological factors underlie the dysfunction, the normal erections from sleep confirming healthy vascular and neurological function. Most cases of ED are multifactorial in etiology and all markedly lessen quality of life and a person's well-being and can lead to depression and low self-esteem as well as emotional and social isolation. Delayed or absent ejaculation can result from nerve damage in conditions such as diabetes, Parkinson's disease, spinal cord injuries, multiple sclerosis, complications after regions, mainly the glands. In men, the bulbospongiosus muscles have two additional functions. They facilitate emptying of the bulbous part of the penile urethra following urination, micturition. Their reflex contraction during ejaculation is responsible for the pulsatile emission of semen from the penis. Prevertebral plexus and are then distributed to target tissues. Semen is formed as luminal contents from the duct's epididymis, ductus deferens, ampulla of the ductus deferens, and glans prostate. Seminal vesicles are moved into the urethra at the base of the penis by the contraction of smooth muscle in the walls of the structures. Pulsatile emission of semen from the penis is generated by the reflex contraction of the bulbospongiosus muscle that forces semen from the base of the penis and out of the external urethral meatus. Bulbospongiosus muscle is innervated by somatic motor fibers carried in the pudendal nerves 2s4, contraction of the internal urethral sphincter, and periurethral smooth muscle, innervated by the sympathetic part of the visceral nervous system, prevents retrograde ejaculation into the bladder. Major pelvic surgeries and pelvic irradiation. Ejaculation is absent after radical prostatectomy for prostate cancer, which also removes the seminal vesicles, but orgasm is still possible as the pudendal nerve is spared. SSRIs, neuroleptics, alcohol, and recreational drugs. Marijuana, cocaine, and heroin often delay orgasm and therefore ejaculation. As in health, the two coincide, even though the nerves involved are different. Because erectile tissues in the clitoris have similar innervation and blood supply to the penis, vulvar swelling is likely compromised by the same conditions that cause ED in men. However, it appears that this is a rare cause of female sexual dysfunction. Reduced clitoral swelling is rarely symptomatic. Note that phosphodiesterase type 5, PDE5 inhibitors, sildenafil, do not improve female sexual dysfunction, even in conditions such as diabetes. Research confirms that otherwise healthy women with complaints of low sexual arousal have a physiologically normal increase in genital congestion in response to visual sexual stimuli, even though they do not find the stimuli mentally sexually arousing. Loss of genital sexual sensitivity from somatic nerve damage, from multiple sclerosis or diabetes, can be highly symptomatic and preclude orgasm. Medications preventing orgasm in men can also affect women. Superficial transverse perineal muscles. The paired superficial transverse perineal muscles follow a course parallel to the posterior margin of the inferior surface of the perineal membrane, Fig. 572. These flat band-shaped muscles, which are attached to ischial tuberosities and rami, extend medially to the perineal body in the midline and stabilize the perineal body. Superficial features of the external genitalia in women. In women, the clitoris and vestibular apparatus, together with a number of skin and tissue folds, form the vulva, Fig. 573. On either side of the midline are two thin folds of skin termed the labia minora, the region enclosed between them and into which the urethra and vagina open is the vestibule. Anteriorly, the labia minora each bifurcate, forming a medial and a lateral fold. The medial folds unite to form the frenulum of the clitoris that joins the glans clitoris. The lateral folds unite ventrally over the glans clitoris and the body of the clitoris to form the prepuce of the clitoris hood. The body of the clitoris extends anteriorly from the glans clitoris and is palpable deep to the prepuce and related skin. Posterior to the vestibule, the labia minora unite, forming a small transverse fold, the frenulum of the labia minora, the fourchette. Within the vestibule, the vaginal orifice is surrounded to varying degrees by a ring-like fold of membrane, the hymen, which may have a small central perforation or may completely close the vaginal opening. Following rupture of the hymen resulting from first sexual intercourse or injury, irregular remnants of the hymen fringe the vaginal opening. The orifices of the urethra and the vagina are associated with the openings of glands, the ducts of the periurethral. Glanskeen's glands open into the vestibule, one on each side of the lateral margin of the urethra. The ducts of the greater vestibular glands, Bartholin's glands, open adjacent to the posterolateral margin of the vaginal opening in the crease between the vaginal orifice and remnants of the hymen. Lateral to the labia minora are two broad folds, the labia majora, which unite anteriorly to form the mons pubis. The mons pubis overlies the inferior aspect of the pubic symphysis and is anterior to the vestibule and the clitoris. Posteriorly, the labia majora do not unite and are separated by a depression termed the posterior commissure, which overlies the position of the perineal body in men. Superficial components of the genital organs in men consist of the scrotum and the penis, figure 5.74. The scrotum is the male homologue of the labia majora in women. In the fetus, labioscrotal swellings fuse across the midline, resulting in a single scrotum into which the testes, figure 5.74, superficial features of the perineum in men. A. Overview. B. Close-up of external genitalia, 506, and their associated musculofascial coverings, blood vessels, nerves, lymphatics, and drainage ducts descend from the abdomen. The remnant of the line of fusion between the labioscrotal swellings and the fetus is visible on the skin of the scrotum as a longitudinal midline raphe that extends from the anus over the scrotal sac and onto the inferior aspect of the body of the penis. The penis consists of a root and body. The attached root of the penis is palpable posterior to the scrotum in the urogenital triangle of the perineum. The pendulous part of the penis body of penis is entirely covered by skin. The tip of the body is covered by the glans penis. The external urethral orifice is a sagittal slit, normally positioned at the tip of the glans. The inferior margin of the urethral orifice is continuous with a midline raphe of the penis, which represents a line of fusion formed in the glans as the urethra develops in the fetus. The base of this raphe is continuous with the frenulum of the glans, which is a median fold of skin that attaches the glans to more loosely attached skin proximal to the glans. The base of the glans is expanded to form a raised circular margin, the corona of the glans. The two lateral ends of the corona join inferiorly at the midline raphe of the glans. The depression posterior to the corona is the neck of the glans. Normally, a fold of skin at the neck of the glans is continuous anteriorly with thin skin that tightly adheres to the glans and posteriorly with thicker skin loosely attached to the body. This fold, known as the prepuce, extends forward to cover the glans. The prepuce is removed during male circumcision, leaving the glans exposed. Superficial fascia of the urogenital triangle. The superficial fascia of the urogenital triangle is continuous with similar fascia on the anterior abdominal wall. As with the superficial fascia of the abdominal wall, the perineal fascia has a membranous layer on its deep surface. This membranous layer Cole's fascia is attached and posteriorly to the perineal membrane, and therefore does not extend into the anal triangle, figure 5.75, and to the ischiopubic rami that form the lateral borders of the urogenital triangle, and therefore does not extend into the thigh, figure 5.5. It defines the external limits of the superficial perineal pouch, lines the scrotum or labia, and extends around the body of the penis and clitoris. Anteriorly, the membranous layer of fascia is continuous over the pubic symphysis and pubic bones, with the membranous layer of fascia on the anterior abdominal wall. In the lower lateral abdominal wall, the membranous layer of abdominal fascia is attached to the deep fascia of the thigh, just inferior to the inguinal ligament, because the membranous layer of fascia encloses the superficial perineal pouch and continues up the anterior abdominal wall. Fluids or infectious materials that accumulate in the pouch can track out of the perineum and onto the lower abdominal wall. This material will not track into the anal triangle or the thigh because the fascia fuses with deep tissues at the borders of these regions. In the clinic, urethral rupture. Urethral rupture may occur at a series of well-defined anatomical points. The commonest injury is a rupture of the proximal spongy urethra below the perineal membrane. The urethra is usually torn when structures of the perineum are caught between a hard object, e.g. a steel beam or crossbar of a bicycle, and the inferior pubic arch. Urine escapes through the rupture into the superficial perineal pouch and descends into the scrotum and up onto the anterior abdominal wall deep to the superficial fascia. In association with severe pelvic fractures, urethral rupture may occur at the prostatomembranous junction above the deep perineal pouch. The urine will extravasate into the true pelvis. The worst and most serious urethral rupture is related to serious pelvic injuries where there is complete disruption of the puboprostatic ligaments. The prostate is dislocated superiorly not only by the ligamentous disruption, but also by the extensive hematoma formed within the true pelvis. The diagnosis can be made by palpating the elevated prostate during a digital rectal examination. Somatic nerves, pudendal nerve. The major somatic nerve of the perineum is the pudendal nerve. This nerve originates from the sacral plexus and carries fibers from spinal cord levels S2 to S4. It leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle, passes around the sacrospinous ligament, and then enters the anal triangle of the perineum by passing medially through the lesser sciatic foramen. As it enters and courses through the perineum, it travels along the lateral wall of the ischio-anal fossa in the pudendal canal, which is a tubular compartment formed in the fascia that covers the obturator internus muscle. This pudendal canal also contains the internal pudendal artery and accompanying veins. The pudendal nerve, figure 5.76, has three major terminal branches: the inferior rectal and perineal nerves and the dorsal nerve of the penis or clitoris, which are fig 5.76, pudendal nerve, A in men, accompanied by branches of the internal pudendal artery, fig 5.20. The inferior rectal nerve is often multiple, penetrates through the fascia of the pudendal canal, and courses medially across the ischio-anal fossa to innervate the external anal sphincter and related regions of the levator ani muscles. The nerve is also general sensory for the skin of the anal triangle and the perineal nerve passes into the urogenital triangle and gives rise to motor and cutaneous branches. The motor branches supply skeletal muscles in the superficial and deep perineal pouches. The largest of the sensory branches is the posterior scrotal nerve in men and the posterior labial nerve in women. The dorsal nerve of the penis and clitoris enters the deep perineal pouch, figure 576. It passes along the lateral margin of the pouch and then exits by passing inferiorly through the perineal membrane in a position just inferior to the pubic symphysis where it meets the body of the clitoris or the penis. It courses along the dorsal surface of the body to reach the glands. The dorsal nerve is sensory to the penis and clitoris, particularly to the glands. Other somatic nerves that enter the perineum are mainly sensory and include branches of the ilioinguinal, genitofemoral, posterior femoral cutaneous, and anococcygeal nerves. Visceral nerves enter the perineum by two routes, and those to the skin, which consist mainly of postganglionic sympathetics, are delivered into the region along the pudendal nerve. These fibers join the pudendal nerve from gray rami communicantes that connect pelvic parts of the sympathetic trunks to the anterior rami of the sacrospinal nerves, CP 481 and figure 5.62. The nose to erectile tissues enter the region mainly by passing through the deep perineal pouch from the inferior hypogastric plexus in the pelvic cavity, CP 488 and Fig 5.63b. The fibers that stimulate erection are parasympathetic fibers, which enter the inferior hypogastric plexus via pelvic splanchnic nerves from spinal cord levels of S2 to S4, see figure 5.63ab. Blood vessels, arteries. The most significant artery of the perineum is the internal pudendal artery, figure 5.77. Other arteries entering the area include the external pudendal, the testicular, and the cremasteric arteries. Internal pudendal artery. The internal pudendal artery originates as a branch of the anterior trunk of the internal iliac artery in the pelvis, figure 5.77. Along with the pudendal nerve, it leaves the pelvis through the greater sciatic foramen inferior to the piriformis muscle. It passes around the ischiospine where the artery lies lateral to the nerve, enters the perineum by coursing through the lesser sciatic foramen, and accompanies the pudendal nerve in the pudendal canal on the lateral wall of the ischio-anal fossa. The branches of the internal pudendal artery are similar to those of the pudendal nerve in the perineum and include the inferior, rectal and perineal arteries, and branches to the erectile tissues of the penis and clitoris, figure 577. Inferior rectal arteries. One or more inferior rectal arteries originate from the internal pudendal artery in the anal triangle and cross the ischio-anal fossa medially to branch and supply muscle and related skin, fig 5.5. They anastomose with middle and superior rectal arteries from the internal iliac artery and the inferior mesenteric artery, respectively, to form a network of vessels that supply the rectum and anal canal. Perineal artery. The perineal artery originates near the anterior end of the pudendal canal and gives off a transverse perineal branch and a posterior scrotal or labial artery to surrounding tissues and skin, figure 5. And terminal part of the internal pudendal artery. The terminal part of the internal pudendal artery accompanies the dorsal nerve of the penis or clitoris into the deep perineal pouch and supplies branches to the tissues in the deep perineal pouch and erectile tissues. Branches that supply the erectile tissues in men include the artery to the bulb of the penis, the urethral artery, the deep artery of the penis, and the dorsal artery of the penis, fig 577. The artery of the bulb of the penis has a branch that supplies the bulbourethral gland and then penetrates the perineal membrane to supply the corpus spongiosum. A urethral artery also penetrates the perineal membrane and supplies the penile urethra and surrounding erectile tissue to the glands. Near the anterior margin of the deep perineal pouch, The internal pudendal artery bifurcates into two terminal branches. A deep artery of the penis penetrates the perineal membrane to enter the crus and supply the crus and corpus cavernosum of the body. The dorsal artery of the penis penetrates the anterior margin of the perineal membrane to meet the dorsal surface of the body of the penis. The vessel courses along the dorsal surface of the penis, medial to the dorsal nerve, and supplies the glans penis and superficial tissues of the penis. It also anastomoses with branches of the deep artery of the penis and the urethral artery. Branches that supply the erectile tissues in women are similar to those in men. And arteries of the bulb of the vestibule supply the bulb of the vestibule and related vagina. Deep arteries of the clitoris supply the crura and corpus cavernosum of the body, and dorsal arteries of the clitoris supply surrounding tissues in the glands. External pudendal arteries. The external pudendal arteries consist of a superficial vessel and a deep vessel, which originate from the femoral artery in the thigh. They course medially to enter the perineum anteriorly and supply related skin of the penis and scrotum, or the clitoris and labia majora. Testicular and cremasteric arteries. In men, the testicular arteries originate from the abdominal aorta and descend into the scrotum through the inguinal canal to supply the testes. Also, cremasteric arteries, which originate from the inferior epigastric branch of the external iliac artery, accompany the spermatic cord into the scrotum. In women, small cremasteric arteries follow the round ligament of the uterus through the inguinal canal. Veins. Veins in the perineum generally accompany the arteries and join the internal pudendal veins that connect with the internal iliac vein in the pelvis, figure 5.578. The exception is the deep dorsal vein of the penis or clitoris that drains mainly the glands and the corpora cavernosa. The deep dorsal vein courses along the midline between the figure 5.78 perineal veins, dorsal arteries on each side of the body of the penis or clitoris, passes through the gap between the inferior pubic ligament and the deep perineal pouch, and connects with the plexus of veins surrounding the prostate in men or bladder in women. External pudendal veins, which drain anterior parts of the labia majora or the scrotum and overlap with the area of drainage of the internal pudendal veins, connect with the femoral vein in the thigh. Superficial dorsal veins of the penis or clitoris that drain skin are tributaries of the external pudendal veins. Lymphatics. Lymphatic vessels from deep parts of the perineum accompany the internal pudendal blood vessels and drain mainly into internal iliac nodes in the pelvis. Lymphatic channels from superficial tissues of the penis or the clitoris accompany the superficial external pudendal blood vessels and drain mainly into superficial inguinal nodes, as do lymphatic channels from the scrotum or labia majora, figure 5.79. The glans penis, glans clitoris, labia minora, and terminal inferior end of the vagina drain into deep inguinal nodes and external iliac nodes. Lymphatics from the testes drain via channels that ascend in the spermatic cord, pass through the inguinal canal, and course up the posterior abdominal wall to connect directly with lateral aortic or lumbar nodes and pre-aortic nodes around the aorta at approximately vertebral levels, Lee and Lei. Therefore, disease from the testes tracks superiorly to nodes high in the posterior abdominal wall and not to inguinal or iliac nodes. Surface anatomy of the pelvis and perineum. Palpable bony features of landmarks for the pelvis are used as locating soft tissue structures, and visualizing the orientation of the pelvic inlet and defining the margins of the perineum. The ability to recognize the normal appearance of structures in the perineum is an essential part of a physical examination. In women, the cervix can be visualized directly by opening the vaginal canal using a speculum. In men, the size and texture of the prostate and the pelvic cavity can be assessed by digital palpation through the anal aperture. Orientation of the pelvis and perineum in the anatomical position. In the anatomical position, the anterior superior iliac spines and the anterior superior edge of the pubic symphysis lie in the same vertical plane. The pelvic inlet faces anterosuperiorly. The urogenital triangle of the perineum is oriented in an almost horizontal plane and faces inferiorly, whereas the anal triangle is more vertical and faces posteriorly. Figs 5.8 over 5.81. How to define the margins of the perineum. The pubic symphysis, ischial tuberosities, and tip of the sacrum are palpable on patients and can be used to define the boundaries of the perineum. This is best done with patients lying on their backs, with their thighs flexed and abducted in the lithotomy position. Fig 582. The ischial tuberosities are palpable on each side as large bony masses near the crease of skin, gluteal fold, between the thigh and gluteal region. They mark the lateral corners of the diamond-shaped perineum. The tip of the coccyx is palpable in the midline posterior to the anal aperture and marks the most posterior limit of the perineum. The anterior limit of the perineum is the pubic symphysis. In women, this is palpable in the midline deep to the foot. Figure 5.8000 lateral view of the pelvic area with the position of the skeletal features indicated. The orientation of the pelvic inlet, urogenital triangle, and anal triangle is also shown. A in a woman, B in a man. Figure 5.8, one anterior view of the pelvic area. A in a woman showing the position of the pubic symphysis. B in a man showing the position of the pubic tubercle, pubic symphysis, and anterior superior iliac spine. Figure 5.82b in a woman, mons pubis. In men, the pubic symphysis is palpable immediately superior to where the body of the penis joins the lower abdominal wall. Imaginary lines that join the ischial tuberosities with the pubic symphysis in front and with the tip of the coccyx behind outline the diamond-shaped perineum. An additional line between the ischial tuberosities divides the perineum into two triangles, the urogenital triangle anteriorly and anal triangle posteriorly. This line also approximates the position of the posterior margin of the perineal membrane. The midpoint of this line marks the location of the perineal body or central tendon of the perineum. Identification of structures in the anal triangle. The anal triangle is the posterior half of the perineum. The base of the triangle faces anteriorly and is an imaginary line joining the two ischial tuberosities. The apex of the triangle is the tip of the coccyx. The lateral margins can be approximated by lines joining the coccyx to the ischial tuberosities. In both women and men, the major feature of the anal triangle is the anal aperture in the center of the triangle. Fat fills the ischioanal fossa on each side of the anal aperture. Figure 5.83. Figure 5 anal triangle with the anal aperture indicated. A in a man, B in a woman. Identification of structures in the urogenital triangle of women. The urogenital triangle is the anterior half of the perineum. The base of the triangle faces posteriorly and is an imaginary line joining the two ischial tuberosities. The apex of the triangle is the pubic symphysis. The lateral margins can be approximated by lines joining the pubic symphysis to the ischial tuberosities. These lines overlie the ischiopubic rami, which can be felt on deep palpation. In women, the major contents of the urogenital triangle are the clitoris, the vestibule, and skin folds that together form the vulva. Figure 5.8 4AB. Two thin skin folds, the labia minora, enclose between them a space termed the vestibule, into which the vagina and the urethra open. Figure 5.84c. Gentle lateral traction on the labia minora opens the vestibule and reveals a soft tissue mound on which the urethra opens. The pararethral skenes glands, one on each side, open into the skin crease between the urethra and the labia minora. Fig 5.84d. Posterior to the urethra is the vaginal opening. The vaginal opening introitus is ringed by remnants of the hymen that originally closes the vaginal orifice and is usually ruptured during the first sexual intercourse. The ducts of the greater vestibular Bartholin's glands, one on Fig. 5.84 structures in the urogenital triangle of a woman. A. Inferior view of the urogenital triangle of a woman with major features indicated. B. Inferior view of the vestibule. The labia minora have been pulled apart to open the vestibule. Also indicated are the glans clitoris, the clitoral hood, and the frenulum of the clitoris. C. Inferior view of the vestibule showing the urethral and vaginal orifices and the hymen. The labia minora have been pulled further apart than in figure 5.84b. D. Inferior view of the vestibule with the left labium minus pulled to the side to show the regions of the vestibule into which the greater vestibular and periurethral glands open. Fig. 5.84 Conti. View through the vaginal canal of the cervix. F. Inferior view of the urogenital triangle of a woman with the erectile tissues of the clitoris and vestibule and the greater vestibular glands indicated with overlays, each side open into the skin crease between the hymen and the adjacent labium minus figure 5.84d. The labia minora each bifurcate anteriorly into medial and lateral folds. The medial folds unite at the midline to form the frenulum of the clitoris. The larger lateral folds also unite across the midline to form the clitoral hood or prepuce that covers the glans clitoris and distal parts of the body of the clitoris. Posterior to the vaginal orifice, the labia minora join, forming a transverse skin fold. The fourchette. The labia majora are broad folds positioned lateral to the labia minora. They come together in front to form the mons pubis, which overlies the inferior aspect of the pubic symphysis. The posterior ends of the labia majora are separated by a depression termed the posterior commissure, which overlies the position of the perineal body. The cervix is visible when the vaginal canal is opened with a speculum, figure 5.84e. The external cervical OS opens onto the surface of the dome-shaped cervix. A recess or gutter, termed the fornix, occurs between the cervix and the vaginal wall and is further subdivided based on location into anterior, posterior, and lateral fornices. The roots of the clitoris occur deep to surface features of the perineum and are attached to the ischiopubic rami and the perineal membrane. The bulbs of the vestibule, figure 5.84f, composed of erectile tissues, lie deep to the labia minora on either side of the vestibule. These erectile masses are continuous via thin bands of erectile tissues with the glans clitoris, which is visible under the clitoral hood. The greater vestibular glands occur posterior to the bulbs of the vestibule on either side of the vaginal orifice. The crura of the clitoris are attached, one on each side, to the ischiopubic rami. Each crus is formed by the attached part of the corpus cavernosum. Interiorly, these erectile corpora detach from bone, curve postero-inferiorly, and unite to form the body of the clitoris. The body of the clitoris underlies the ridge of skin immediately anterior to the clitoral hood. Prepuce, the glans clitoris is positioned at the end of the body of the clitoris. Identification of structures in the urogenital triangle of men. In men, the urogenital triangle contains the root of the penis. The testes and associated structures, although they migrate into the scrotum from the abdomen, are generally evaluated with the penis during a physical examination. The scrotum in men is homologous to the labia majora in women. Each oval testis is readily palpable through the skin of the scrotum, figure 5.85a. Posterolateral to the testis is an elongated mass of tissue, often visible as a raised ridge that contains lymphatics and blood vessels of the testis, and the epididymis and ductus deferens. A midline raphe, figure 5.85b, is visible on the skin separating left and right sides of the scrotum. In some individuals, this raphe is prominent and extends from the anal aperture over the scrotum and along the ventral surface of the body of the penis to the frenulum of the glans. The root of the penis is formed by the attached parts of the corpus spongiosum and the corpora cavernosa. The corpus spongiosum is attached to the perineal membrane and can be easily palpated as a large mass anterior to the perineal body. This mass, which is covered by the bulbal spongiosus muscles, is the bulb of penis. The corpus spongiosum detaches from the perineal membrane anteriorly, becomes the ventral part of the body of the penis shaft of penis, and eventually terminates as the expanded glans penis figure 5.8 5CD. The crura of the penis, one crus on each side, are the attached parts of the corpora cavernosa and are anchored to the ischiopubic rami figure 5.8 5E. The corpora cavernosa are unattached anteriorly and come the paired erectile masses that form the dorsal part of the body of the penis. The glans penis caps the anterior ends of the corpora cavernosa, figure 5.8. 5 structures in the urogenital triangle of a man. A. Inferior view. B. Ventral surface of the body of the penis. 520. Figure 5.85. Con C. Anterior view of the glans penis showing the urethral opening. D. Lateral view of the body of the penis and glans. E. Inferior view of the urogenital triangle of a man with the erectile tissues of the penis indicated with overlays. Clinical cases. Case 1. Varicocele. A 25-year-old man visited his family physician because he had a dragging feeling in the left side of his scrotum. He was otherwise healthy and had no other symptoms. During examination, the physician palpated the left testis, which was normal, although he noted soft nodular swelling around the superior aspect of the testes and the epididymis. In his clinical notes, he described these findings as a bag of worms, figure 5.86. The bag of worms was a varicocele. The venous drainage of the testis is via the pampiniform plexus of veins that runs within the spermatic cord. A varicocele is a collection of dilated veins that arise from the pampiniform plexus. In many ways, they are similar to varicose veins that develop in the legs. Typically, the patient complains of a dragging feeling in the scrotum and around the testis, which is usually worse toward the end of the day. The family physician recommended surgical treatment, with a recommendation for surgery through an inguinal incision. A simple surgical technique divides the skin around the inguinal ligament. The aponeurosis of the external oblique muscle is divided in the anterior abdominal wall to display the spermatic cord. Careful inspection of the spermatic cord reveals the veins, which are surgically ligated. Another option is to embolize the varicocele. In this technique, a small catheter is placed via the right femoral vein. The catheter is advanced along the external iliac vein and the common iliac vein and into the inferior vena cava. The catheter is then positioned in the left renal vein, and a venogram is performed to demonstrate the origin of the left testicular vein. The catheter is advanced down the left testicular vein into the veins of the inguinal canal and the pampiniform plexus. Metal coils to occlude the vessels are injected, and the catheter is withdrawn. The patient asked how blood would drain from the testis after the operation. Although the major veins of the testis had been occluded, small collateral veins running within the scrotum and around the outer aspect of the spermatic cord permitted drainage without recurrence of the varicocele. Figure 5.86 left testicular venogram demonstrating the pampiniform plexus of veins. Case 2, pelvic kidney. A young woman visited her family practitioner because she had mild upper abdominal pain. An ultrasound demonstrated gallstones within the gallbladder, which explained the patient's pain. However, when the technician assessed the pelvis, she noted a mass behind the bladder, which had sonographic findings similar to a kidney, figure 5.87. What did the sonographer do next? Having demonstrated this pelvic mass behind the bladder, the sonographer assessed both kidneys. The patient had a normal right kidney. However, the left kidney could not be found in its usual place. The technician diagnosed a pelvic kidney. A pelvic kidney can be explained by the embryology. The kidneys develop from a complex series of structures that originate adjacent to the bladder within the fetal pelvis. As development proceeds, and the functions of the various parts of the developing kidneys change, they attain a superior position in the upper abdomen, adjacent to the abdominal aorta and inferior vena cava, on the posterior abdominal wall. A developmental arrest or complication may prevent the kidney from obtaining its usual position. Fortunately, it is unusual for patients to have any symptoms relating to a pelvic kidney. This patient had no symptoms attributable to the pelvic kidney, and she was discharged. Fig. 5.87 Sagittal computed tomogram demonstrating a pelvic kidney. Case 3. Ovarian torsion. A 19-year-old woman presented to the emergency department with a 36-hour history of lower abdominal pain that was sharp and initially intermittent, later becoming constant and severe. The patient also reported feeling nauseated and vomited once in the ER. She did not have diarrhea and had opened her bowels normally 8 hours before admission. She had no symptoms of dysuria. She was afebrile, slightly tachycardic at 95 min, and had a normal blood pressure. Blood results showed mild leukocytosis of 11.6x109 and normal renal and liver function tests. She reported being sexually active with a long-term partner. She was never pregnant, and the urine pregnancy test on admission was negative. On physical examination, there was tenderness in the right iliac fossa with guarding. On vaginal examination, a tender mass in the right adnexal region was felt. The patient subsequently underwent a transvaginal ultrasound examination for evaluation of adnexal pathology. The scan showed a markedly enlarged right ovary, measuring up to 8 centimeters in long axis with echogenic stroma and peripherally distributed follicles. There was no internal vascularity when color Doppler was applied. A small amount of free fluid was seen in the pouch of Douglas. The diagnosis of ovarian torsion was made. Ovarian torsion is the twisting of an ovary on its suspensory ligament, which contains arterial, venous, and lymphatic vessels, forming so-called vascular pedicle, leading to a compromised blood supply. Initially, the venous and lymphatic circulation is compromised, resulting in ovarian edema and enlargement. The arterial flow is maintained longer due to thicker and less compressible arterial walls. Prolonged torsion leads to increased internal ovarian pressure that eventually results in arterial thrombosis, ischemia of the ovarian tissue, and necrosis. If the correct diagnosis and treatment are delayed, the patient may develop generalized sepsis. The symptoms are nonspecific, making the diagnosis of ovarian torsion challenging. There is often no significant past medical history. At surgery, the right ovary was hemorrhagic and necrotic, with the pedicle twisted 360 degrees. The left ovary was normal in appearance. Right-sided salpingo-oophorectomy was performed, and histopathological examination confirmed completely necrotic ovary without any residual normal ovarian tissue. The patient made a quick recovery after surgical intervention. Ovarian torsion is encountered in women of all ages, but those of reproductive age have much higher prevalence. Torsion of a normal ovary is uncommon and is seen more frequently in adolescent population, with elongated pelvic ligaments, fallopian tube spasm, or more mobile fallopian tubes or mesosalpinx cited as contributing factors. Case 4. Sciatic nerve compression. A young man developed pain in his right gluteal region in the posterior aspect of the thigh and around the posterior and lateral aspects of the leg. On further questioning, he reported that the pain also radiated over the lateral part of the foot, particularly around the lateral malleolus. The areas of pain correspond to dermatomes L4 to S3 nerves. Over the following weeks, the patient began to develop muscular weakness, predominantly foot drop. These findings are consistent with loss of the motor function and sensory change in the common fibular nerve, which is a branch of the sciatic nerve in the lower limb. A computed tomography CT scan of the abdomen and pelvis revealed a mass in the posterior aspect of the right side of the pelvis. The mass was anterior to the piriformis muscle and adjacent to the rectum. On the anterior belly of the piriformis muscle, the sciatic nerve is formed from the roots of L4 to S3 nerves. The mass in the patient's pelvis compressed this nerve, producing his sensory and motor dysfunction. During surgery, the mass was found to be a benign nerve tumor and was excised. This patient had no long-standing neurological deficit. Case 5. Left common iliac artery obstruction. A 65-year-old man was examined by a surgical intern because he had a history of buttock pain and impotence. On examination, he had a reduced peripheral pulse on the left foot compared to the right. On direct questioning, the patient revealed that he experienced severe left-sided buttock pain after walking 100 yards. After a short period of rest, he could walk another 100 yards before the same symptoms recurred. He also noticed that over the past year, he was unable to obtain an erection. He smoked heavily and was on no other drugs or treatment. The pain in the left buttock is ischemic in nature. He gives a typical history relating to lack of blood flow to the muscles. A similar finding is present when muscular branches of the femoral artery are occluded or stenosed. Such patients develop similar ischemic pain in the calf muscles called intermittent claudication. How does the blood get to the gluteal muscles? Blood arrives at the aortic bifurcation and then passes into the common iliac arteries, which divide into the internal and external iliac vessels. The internal iliac artery then divides into anterior and posterior divisions, which in turn give rise to vessels that leave the pelvis by passing through the greater sciatic foramen and supply the gluteal muscles. The internal pudendal artery also arises from the anterior division of the internal iliac artery and supplies the penis. The patient's symptoms occur on the left side, suggesting that an obstruction exists on that side only. Because the patient's symptoms occur on the left side only, the lesion is likely in the left common iliac artery efig 5 flow and is preventing blood flow into the external and internal iliac arteries on the left side. Continues. Case 5. Cond. How will I be treated? Asked the patient. The patient was asked to stop smoking and begin regular exercise. Other treatment options include unblocking the lesion by ballooning the blockage to reopen the vessels or by a surgical bypass graft. Stopping smoking and regular exercise improved the patient's walking distance. The patient underwent the less invasive procedure of ballooning the vessel angioplasty, and as a result, he was able to walk unhindered and to have an erection. Case 6. Iatrogenic ureteric injury. A 50-year-old woman was admitted to hospital for surgical resection of the uterus hysterectomy for cancer. The surgeon was also going to remove all the pelvic lymph nodes and carry out a bilateral salpingo-oophorectomy, removal of uterine tubes and ovaries. The patient was prepared for this procedure and underwent routine surgery. 25 hours after surgery, it was noted that the patient had passed no urine and her abdomen was expanding. An ultrasound scan demonstrated a considerable amount of fluid within the abdomen. Fluid withdrawn from the abdomen was tested and found to be urine. It was postulated that this patient's ureters had been damaged during the surgery. The pelvic part of the ureter courses postero-inferiorly and external to the parietal peritoneum on the lateral wall of the pelvis anterior to the internal iliac artery. It continues in its course to a point approximately 2 cm superior to the ischial spine, and then passes anteromedially and superior to the levator ani muscles. Importantly, the ureter closely adheres to the peritoneum. The only structure that passes between the ureter and the peritoneum in men is the ductus deferens. In women, however, as the ureter descends on the pelvic wall, it passes under the uterine artery. The ureter continues close to the lateral fornix of the vagina, especially on the left, and enters the posterior-superior angle of the bladder. It was at this point that the ureter was inadvertently damaged. Ectopic pregnancy. A 25-year-old woman was admitted to the emergency department with a complaint of pain in her right iliac fossa. The pain had developed rapidly over approximately 40 minutes and was associated with cramps and vomiting. The surgical intern made an initial diagnosis of appendicitis. The typical history for appendicitis is a central abdominal, colicky, intermittent waxing and waning pain, which over a period of hours localizes to become a constant pain in the right iliac fossa. The central colicky pain is typical for a poorly localized visceral type of pain. As the parietal peritoneum becomes inflamed, the pain becomes localized. Although this patient does have right iliac fossa pain, the history is not typical for appendicitis, although it must be remembered that patients may not always have a classical history for appendicitis. The surgical intern asked a more senior colleague for an opinion. The senior colleague considered other anatomical structures that lie within the right iliac fossa as a potential cause of pain. These include the appendix, the cecum, and the small. Case 7. Knowing the anatomy and recognizing the possibility of ureteric damage enabled the surgeons to reestablish continuity of the ureter surgically. The patient was hospitalized a few days longer than expected and made an uneventful recovery. Bowel, musculoskeletal pain and referred pain could also be potential causes. In women, pain may also arise from the ovary, fallopian tube, and uterus. In a young patient, diseases of these organs are rare. Infection and pelvic inflammatory disease may occur in the younger patient and need to be considered. The patient gave no history of these disorders. Upon further questioning, however, the patient revealed that her last menstrual period was 6 weeks before this examination. The senior physician realized that a potential cause of the abdominal pain was a pregnancy outside the uterus, ectopic pregnancy. The patient was rushed for an abdominal ultrasound, which revealed no fetus or sac in the uterus. She was also noted to have a positive pregnancy test. The patient underwent surgery and was found to have a ruptured fallopian tube caused by an ectopic pregnancy. Whenever a patient has apparent pelvic pain, it is important to consider the gender-related anatomical differences. Ectopic pregnancy should always be considered in women of childbearing age. Case 8. Uterine tumor. A 35-year-old woman visited her family practitioner because she had a bloating feeling and an increase in abdominal girth. The family practitioner examined the lower abdomen, which revealed a mass that extended from the superior pubic rami to the level of the umbilicus. The superior margin of the mass was easily palpated, but the inferior margin appeared to be less well defined. This patient has a pelvic mass. When examining a patient in the supine position, the observer should uncover the whole of the abdomen. Inspection revealed a bulge in the lower abdomen to the level of the umbilicus. Palpation revealed a hard and slightly irregular mass with well-defined superior and lateral borders and a less well-defined inferior border, giving the impression that the mass continued into the pelvis. The lesion was dull to percussion. Auscultation did not reveal any abnormal sounds. The doctor pondered which structures this mass may be arising from. When examining the pelvis, it is important to remember the sex differences. Common to both men and women are the rectum, bowel, bladder, and musculature. Certain pathological states are also common to both sexes, including the development of pelvic abscesses and fluid collections. In men, the prostate cannot be palpated transabdominally, and it is extremely rare for it to enlarge to such an extent in benign diseases. Aggressive prostate cancer can spread throughout the whole of the pelvis, although this is often associated with bowel obstruction and severe bladder symptoms. In women, a number of organs can develop large masses, including the ovaries, solid and cystic tumors, the embryological remnants within the broad ligaments, and the uterus, pregnancy, and fibroids. The physician asked further questions. It is always important to establish whether the patient is pregnant. Occasionally, pregnancy may come as a surprise to the patient. This patient's pregnancy test was negative. After the patient emptied her bladder, there was no change in the mass. The physician thought the mass might be a common benign tumor of the uterus, fibroid. To establish the diagnosis, he obtained an ultrasound scan of the pelvis, which confirmed that the mass stemmed from the uterus. The patient was referred to a gynecologist, and after a long discussion regarding her symptomatology, fertility, and risks, the surgeon and the patient agreed that a hysterectomy, surgical removal of the uterus, would be an appropriate course of therapy. The patient sought a series of opinions from other gynecologists, all of whom agreed that surgery was the appropriate option. The fibroid was removed with no complications. Case 9. Uterine fibroids. A 52-year-old woman was referred to a gynecologist. Magnetic resonance imaging (MRI) indicated the presence of uterine fibroids. After a long discussion regarding her symptomatology, fertility, and risks, she was offered the choice between a hysterectomy, surgical removal of the uterus, or uterine artery embolization. A uterine artery embolization is a procedure where an interventional radiologist uses a catheter to inject small particles into the uterine arteries. This reduces the blood supply to the fibroids and causes them to shrink. The patient opted for the uterine artery embolization. An MRI performed 6 months after the embolization procedure showed a favorable reduction in the size of the uterine fibroids EFIG 5.89. EFIG 5.89 sagittal MRI of the pelvic cavity. A. Measurement of a fibroid before the uterine artery embolization. B. Measurement of a fibroid 6 months after the embolization. The size of the fibroid has decreased. Arteries 653 veins, 655 nerves, 655. Surface anatomy 659. Lower limb. Surface anatomy 659, avoiding the sciatic. Nerve 659, finding the femoral artery in the femoral triangle 660, identifying structures around the knee 660, visualizing the contents of the popliteal fossa 660, 2. Finding the tarsal tunnel, the gateway to the foot 663, identifying tendons around the ankle, and in the foot 664, finding the dorsalis pedis artery 665, approximating the position of the plantar arterial arch, 665 major superficial veins, 666 pulse points, 667 clinical cases, 668 conceptual overview. General introduction. The lower limb is directly anchored to the axial skeleton by a sacroiliac joint and by strong ligaments, which link the pelvic bone to the sacrum. It is separated from the abdomen, back, and perineum by a continuous line, figure 6.1, which joins the pubic tubercle with the anterior superior iliac spine position of the inguinal ligament, and then continues along the iliac crest to the posterior superior iliac spine to separate the lower limb from the anterior and lateral abdominal walls, then passes between the posterior superior iliac spine and along the dorsolateral surface of the sacrum to the coccyx to separate the lower limb from the muscles of the back, and joins the medial margin of the sacrotuberous ligament, the ischial tuberosity, the ischial-pubic ramus, and the pubic symphysis to separate the lower limb from the perineum. The lower limb is divided into the gluteal region, thigh, leg, and foot on the basis of major joints, component bones, and superficial landmarks, Fig. 6-2. The gluteal region is posterolateral and between the iliac crest and the fold of skin gluteal fold that defines the lower limit of the buttocks. Anteriorly, the thigh is between the inguinal ligament and the knee joint. The hip joint is just inferior to the middle third of the inguinal ligament, and the posterior thigh is between the gluteal fold and the knee, and the leg is between the knee and ankle joint, and the foot is distal to the ankle joint. The femoral triangle and popliteal fossa, as well as the posteromedial side of the ankle, are important areas of transition through which structures pass between regions, figure 6.3. The femoral triangle is a pyramid-shaped depression formed by muscles in the proximal regions of the thigh and by the inguinal ligament, which forms the base of the triangle. The major blood supply and one of the nerves of the limb, femoral nerve, enter into the thigh from the abdomen by passing under the inguinal ligament and into the femoral triangle. The popliteal fossa is posterior to the knee joint and is a diamond-shaped region formed by muscles of the thigh and leg. Major vessels and nerves pass between the thigh and leg through the popliteal fossa. Most nerves, vessels, and flexor tendons that pass between the leg and foot pass through a series of canals, collectively termed the tarsal tunnel on the posteromedial side of the ankle. The canals are formed by adjacent bones and a flexor retinaculum, which holds the tendons in position. Function: support the body weight. A major function of the lower limb is to support the weight of the body with minimal expenditure of energy. When standing erect, the center of gravity is anterior to the edge of the C vertebra in the pelvis, figure 6.4. The vertical line through the center of gravity is slightly posterior to the hip joints, anterior to the knee and ankle joints, and directly over the almost circular support base formed by the feet on the ground, and holds the knee and hip joints in extension. The organization of ligaments at the hip and knee joints, together with the shape of the articular surfaces, particularly at the knee, facilitates locking of these joints into position when standing, thereby reducing the muscular energy required to maintain a standing position. Locomotion. A second major function of the lower limbs is to move the body through space. This involves the integration of movements at all joints in the lower limb to position the foot on the ground and to move the body over the foot. Movements at the hip joint are flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction, figure 6.5. The knee and ankle joints are primarily hinge joints. Movements at the knee are mainly flexion and extension, figure 666a. Movements at the ankle are dorsiflexion, movement of the dorsal side of the foot toward the leg, and plantar flexion, figure 6.6b. During walking, many anatomical features of the lower limbs contribute to minimizing fluctuations in the body's center of gravity, and thereby reduce the amount of energy needed to maintain locomotion and produce a smooth, figure 6.5 movements of the hip joint. A. Flexion and extension. B. Abduction and adduction. C. External and internal rotation. D. Circumduction. Fig. 6.6 movements of the knee and ankle. A. Knee flexion and extension. B. Ankle dorsiflexion and plantar flexion. Efficient gait, figure 6.7. They include pelvic tilt in the coronal plane, pelvic rotation in the transverse plane, movement of the knees toward the midline, flexion of the knees, and complex interactions between the hip, knee, and ankle. As a result, during walking, the body's center of gravity normally fluctuates only 5 cm in both vertical and lateral directions. Component parts, bones and joints. The bones of the gluteal region in the thigh are the pelvic bone and the femur fig. The large ball and socket joint between these two bones is the hip joint. The femur is the bone of the thigh. At its distal end, its major weight-bearing articulation is with the tibia, but it also articulates anteriorly with the patella kneecap. The patella is the largest sesamoid bone in the body and is embedded in the quadriceps femoris tendon. The joint between the femur and tibia is the principal articulation of the knee joint, but the joint between the patella and femur shares the same articular cavity. Although the main movements at the knee are flexion and extension, the knee joint also allows the femur to rotate on the tibia. This rotation contributes to locking of the knee when fully extended, particularly when standing. The leg contains 2 bones. The tibia is medial in position, is larger than the laterally positioned fibula, and is the weight-bearing bone. The fibula does not take part in the knee joint and forms only the most lateral part of the ankle joint. Proximally, it forms a small synovial joint, superior tibiofibular joint, with the inferolateral surface of the head of the tibia. The tibia and fibula are linked along their lengths by an interosseous membrane, and at their distal ends by a fibrous inferior tibiofibular joint, and little movement occurs between them. The distal surfaces of the tibia and fibula together form a deep recess. The ankle joint is formed by this recess and part of one of the tarsal bones of the foot talus, which projects into the recess. The ankle is most stable when dorsiflexed. Figure 6.7, some of the determinants of gait. Figure 6.8, bones and joints of the lower limb. The bones of the foot consist of the tarsal bones, the metatarsals, and the phalanges. Figure 6.9. There are 7 tarsal bones, which are organized in 2 rows with an intermediate bone between the 2 rows on the medial side. Inversion and eversion of the foot, or turning the sole of the foot inward and outward respectively, occur at joints between the tarsal bones. The tarsal bones articulate with the metatarsals at tarsum to tarsal joints, which allow only limited sliding movements. Independent movements of the metatarsals are restricted by deep transverse metatarsal ligaments, which effectively link together the distal heads of the bones at the metatarsophalangeal joints. There is a metatarsal for each of the 5 digits, and each digit has 3 phalanges except for the great toe, digit Y, which has only 2. The metatarsophalangeal joints allow flexion, extension, abduction, and adduction of the digits, but the range of movement is more restricted than in the hand. The terphalangeal joints are hinge joints and allow flexion and extension. The bones of the foot are not organized in a single plane so that they lie flat on the ground. Rather, the metatarsals and tarsals form longitudinal and transverse arches, figure 6.0. The longitudinal arch is highest on the medial side of the foot. The arches are flexible in nature and are supported by muscles and ligaments. They absorb and transmit forces during walking and standing. Muscles of the gluteal region consist predominantly of extensors, rotators, and abductors of the hip joint, figure 6.1.1. In addition to moving the thigh on a fixed pelvis, these muscles also control the movement of the pelvis relative to the limb bearing, the body's weight-bearing or stance limb, while the other limb swings forward swing limb during walking. Fig. 6.1. Muscles of the gluteal region. Major flexor muscles of the hip, iliopsoas, psoas major, and iliacus do not originate in the gluteal region or the thigh. Instead, they are attached to the posterior abdominal wall and descend through the gap between the inguinal ligament and pelvic bone to attach to the proximal end of the femur, figure 6.1.2. Muscles in the thigh and leg are separated into 3 compartments by layers of fascia, bones, and ligaments, figure 6.1.3. In the thigh, there are medial adductor, anterior extensor, and posterior flexor compartments, and most muscles in the medial compartment act mainly on the hip joint. The large muscles hamstrings in the posterior compartment act on the hip extension and knee flexion because they attach to both the pelvis and bones of the leg. Muscles in the jointed compartment, quadriceps femoris, predominantly extend the knee. Muscles in the leg are divided into lateral fibular, anterior, and posterior compartments, and muscles in the lateral compartment predominantly invert the foot. And muscles in the anterior compartment dorsiflex the foot and extend the digits. And muscles in the posterior compartment plantarflex the foot and flex the digits. One of the muscles can also flex the knee because it attaches superiorly to the femur. Specific muscles in each of the 3 compartments in the leg also provide dynamic support for the arches of the foot. Muscles found entirely in the foot, intrinsic muscles, modify the forces produced by tendons entering the toes from the leg and provide dynamic support for the longitudinal arches of the foot when walking, particularly when levering the body forward on the stance limb just before toe off. Fig. 6.1. 2 major flexors of the hip. Relationship to other regions. Unlike in the upper limb, where most structures pass between the neck and limb through a single axillary inlet, in the lower limb, there are 4 major entry and exit points between the lower limb and the abdomen, pelvis, and perineum, figure 6.14. These are in the gap between the inguinal ligament and pelvic bone, the greater sciatic foramen, the obturator canal at the top of the obturator foramen, and the lesser sciatic foramen, abdomen. The lower limb communicates directly with the abdomen through a gap between the pelvic bone and the inguinal ligament, fig. 6.6.14. Structures passing through this gap include: in muscles, psoas major, iliacus, and pectinus, on the nerves, femoral and femoral branch of the genitofemoral nerves, and the lateral cutaneous nerve of the thigh, and vessels, femoral artery and vein, and lymphatics, fig. 6.14, apertures of communication between the lower limb and other regions. This gap between the pelvic bone and the inguinal ligament is a weak area in the abdominal wall and often associated with abnormal protrusion of the abdominal cavity and contents into the thigh, femoral hernia. This type of hernia usually occurs where the lymphatic vessels pass through the gap, the femoral canal. Pelvis. Structures within the pelvis communicate with the lower limb through two major apertures. Fig 614. Posteriorly, structures communicate with the gluteal region through the greater sciatic foramen and include a muscle, piriformis, nerves, sciatic, superior and inferior gluteal, and pudendal nerves, and vessels, superior and inferior gluteal arteries and veins, and the internal pudendal artery. The sciatic nerve is the largest peripheral nerve of the body and is the major nerve of the lower limb. Anteriorly, the obturator nerve and vessels pass between the pelvis and thigh through the obturator canal. This canal is formed between bone at the top of the obturator foramen and the obturator membrane, which closes most of the foramen during life. Perineum. Structures pass between the perineum and gluteal region through the lesser sciatic foramen. Fig 6-4. The most important with respect to the lower limb is the tendon of the obturator internus muscle, the nerve and artery of the perineum. The internal pudendal artery and pudendal nerve pass out of the pelvis through the greater sciatic foramen into the gluteal region, and then immediately pass around the ischial spine and sacrospinous ligament and through the lesser sciatic foramen to enter the perineum. Key points. Innervation is by lumbar and sacrospinal nerves. Somatic motor and general sensory innervation of the lower limb is by peripheral nerves emanating from the lumbar and sacral plexuses on the posterior abdominal and pelvic walls. These plexuses are formed by the anterior rami of Lone to L3, and most of L4 lumbar plexus and L4 to S5 sacral plexus. Nerves originating from the lumbar and sacral plexuses and entering the lower limb carry fibers from spinal cord levels Lone to S3 Fig 615. Nerves from lower sacral segments innervate the perineum. Terminal nerves exit the abdomen and pelvis through a number of apertures and foramina and enter the limb. As a consequence of this innervation, lumbar and upper sacral nerves are tested clinically by examining the lower limb. In addition, clinical signs such as pain, pins and needles sensations, paresthesia, and fascicular muscle twitching resulting from any disorder affecting these spinal nerves, e.g., herniated intervertebral disc in the lumbar region, appear in the lower limb. Dermatomes in the lower limb are shown in Figure 616. Regions that can be tested for sensation and are reasonably autonomous have minimal overlap are over the inguinal ligament, L1, lateral side of the thigh, 2, lateral medial side of the thigh, L3, medial side of the great toe, digit 1, lower medial side of digit 2, L5, center little toe, digit V, S1, back of the thigh, S2, and on skin over the gluteal fold. Dermatomes of S4 and S5 are tested in the perineum. Selected joint movements are used to test myotomes. Fig 617, for example. Fig 616, dermatomes of the lower limb. Dots indicate autonomous zones, i.e. with minimal overlap. Inflection of the hip is controlled primarily by L1 and L2. Extension of the knee is controlled mainly by L3 and L4. And knee flexion is controlled mainly by L5 to S2. And plantar flexion of the foot is controlled predominantly by S1 and S2. Induction of the digits is controlled by S2 and S3. In an unconscious patient, both somatic sensory and somatic motor functions of spinal cord levels can be tested using tendon reflexes, and tap on the patellar ligament at the knee tests predominantly L3 and L4. A tendon tap on the calcaneal tendon posterior to the ankle tendon of gastrocnemius and soleus tests S1 and S2. 2. Each of the major muscle groups or compartments in the lower limb is innervated primarily by one or more of the major nerves that originate from the lumbar and sacral plexuses. Fig 618. Large muscles in the gluteal region are innervated by the superior and inferior gluteal nerves. Major nerves of the lower limb colors indicate regions of motor innervation, and most muscles in the anterior compartment of the thigh are innervated by the femoral nerve, except the tensor fasciae latae, which are innervated by the superior gluteal nerve. Most muscles in the medial compartment are innervated mainly by the obturator nerve, except the pectineus, which is innervated by the femoral nerve, and part of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. And most muscles in the posterior compartment of the thigh and the leg and in the sole of the foot are innervated by the tibial part of the sciatic nerve, except the short head of the biceps femoris in the posterior thigh, which is innervated by the common fibular division of the sciatic nerve. The anterior and lateral compartments of the leg and muscles associated with the dorsal surface of the foot are innervated by the common fibular part of the sciatic nerve. In addition to innervating major muscle groups, each of the major peripheral nerves originating from the lumbar and sacral plexuses carries general sensory information from patches of skin, figure 619. Sensation from these areas can be used to test for peripheral nerve lesions. The femoral nerve innervates skin on the anterior thigh, medial side of the leg, and medial side of the ankle. The obturator nerve innervates the medial side of the thigh. The tibial part of the sciatic nerve innervates the lateral side of the ankle and foot. The common fibular nerve innervates the lateral side of the leg and the dorsum of the foot. Nerves related to bone. The common fibular branch of the sciatic nerve curves laterally around the neck of the fibula when passing from the popliteal fossa into the leg, figure 6.20. The nerve can be rolled against bone just distal to the attachment of biceps femoris to the head of the fibula. In this location, the nerve can be damaged by impact injuries, fractures to the bone, or leg casts that are placed too high. Superficial veins. Large veins embedded in the subcutaneous superficial fascia of the lower limb, figure 6.21, often become distended varicose. These vessels can also be used for vascular transplantation. The most important superficial veins are the great and small saphenous veins, which originate from the medial and lateral sides, respectively, of a dorsal venous arch in the foot. The great saphenous vein passes up the medial side of the leg, knee, and thigh to pass through an opening in deep fascia, covering the femoral triangle, and join with the femoral vein. The small saphenous vein passes behind the distal end of the fibula, lateral malleolus, and up the back of the leg to penetrate deep fascia and join the popliteal vein posterior to the knee. Regional anatomy, bony pelvis. The external surfaces of the pelvic bones, sacrum and coccyx, are predominantly the regions of the pelvis associated with the lower limb, although some muscles do originate from the deep or internal surfaces of these bones and from the deep surfaces of the lumbar vertebrae above figure 6.2.2. Each pelvic bone is formed by three bones, ilium, ischium, and pubis, which fuse during childhood. The ilium is superior, and the pubis and ischium are anteroinferior and posteroinferior, respectively. The ilium articulates with the sacrum. The pelvic bone is further anchored to the end of the vertebral column, sacrum and coccyx, by the sacrotuberous and sacrospinous ligaments, which attach to a tuberosity and spine on the ischium. The outer surface of the ilium and the adjacent surfaces of the sacrum, coccyx, and sacrotuberous ligament are associated with the gluteal region of the lower limb and provide extensive muscle attachment. The ischial tuberosity provides attachment for many of the muscles in the posterior compartment of the thigh, and the ischiopubic ramus and body of the pubis are associated mainly with muscles in the medial compartment of the thigh. The head of the femur articulates with the acetabulum on the lateral surface of the pelvic bone. Ilium, the upper fan-shaped part of the ilium, is associated on its inner side with the abdomen and on its outer side with the lower limb. Top of this region is the iliac crest, which, fig. 6.22, external surface of the bony pelvis, lateral view, ends anteriorly as the anterior superior iliac spine and posteriorly as the posterior superior iliac spine. A prominent lateral expansion of the crest just posterior to the anterior superior iliac spine is the tuberculum of the iliac crest. The anterior inferior iliac spine is on the anterior margin of the ilium, and below this, where the ilium fuses with the pubis, is a raised area of bone, the iliopubic eminence. The gluteal surface of the ilium faces posterolaterally and lies below the iliac crest. It is marked by 3 curved lines, inferior, anterior, and posterior gluteal lines, which divide the surface into 4 regions. The inferior gluteal line originates just superior to the anterior inferior iliac spine and curves inferiorly across the bone to end near the posterior margin of the acetabulum. The rectus femoris muscle attaches to the anterior inferior iliac spine and to a roughened patch of bone between the superior margin of the acetabulum and the inferior gluteal line. The anterior gluteal line originates from the lateral margin of the iliac crest between the anterior superior iliac spine and the tuberculum of the iliac crest and arches inferiorly across the ilium to disappear just superior to the upper margin of the greater sciatic foramen. The gluteus minimus muscle originates from between the inferior and anterior gluteal lines. The posterior gluteal line descends almost vertically from the iliac crest to a position near the posterior inferior iliac spine. The gluteus medius muscle attaches to bone between the anterior and posterior gluteal lines, and the gluteus maximus muscle attaches posterior to the posterior gluteal line. Ischiotuberosity. The ischiotuberosity is postero-inferior to the acetabulum and is associated mainly with the hamstring muscles of the posterior thigh, figure 6.23. It is divided into upper and lower areas by a transverse line. The upper area of the ischiotuberosity is oriented vertically and is further subdivided into 2 parts by an oblique line, which descends from medial to lateral across the surface. The more medial part of the upper area is for the attachment of the combined origin of the semitendinosus muscle and the long head of the biceps femoris muscle. The lateral part is for the attachment of the semimembranosus muscle. The lower area of the ischiotuberosity is oriented horizontally and is divided into medial and lateral regions by a ridge of bone. The lateral region provides attachment for part of the adductor magnus muscle. The medial part faces inferiorly and is covered by connective tissue and by a bursa. When sitting, this medial part supports the body weight. The sacrotuberous ligament is attached to a sharp ridge on the medial margin of the ischiotuberosity, ischiopubic ramus, and pubic bone. The external surfaces of the ischiopubic ramus anterior to the ischiotuberosity and the body of the pubis provide attachment for muscles of the medial compartment of the thigh, figure 6.23. These muscles include the adductor longus, adductor brevis, adductor magnus, pectinus, and gracilis. Acetabulum. The large cup-shaped acetabulum, for articulation with the head of the femur, is on the lateral surface of the pelvic bone in the region where the ilium, pubis, and ischium fuse, figure 6.24. The margin of the acetabulum is marked inferiorly by a prominent notch, acetabular notch. The wall of the acetabulum consists of non-articular and articular parts. The non-articular part is rough and forms a shallow circular depression. The acetabular fossa in central and inferior parts of the acetabular floor. The acetabular notch is continuous. The acetabular fossa. The articular surface is broad and surrounds the interior, superior, and posterior margins of the acetabular fossa. The smooth, crescent-shaped articular surface, the lunate surface, is broadest superiorly, where most of the body's weight is transmitted through the pelvis to the femur. The lunate surface is deficient inferiorly at the acetabular notch. The acetabular fossa provides attachment for the ligament of the head of the femur, whereas blood vessels and nerves pass through the acetabular notch. In the clinic, pelvic fractures. The pelvic bone, sacrum, and associated joints form a bony ring surrounding the pelvic cavity. Soft tissue and visceral organ damage must be suspected when the pelvis is fractured. Patients with multiple injuries and evidence of chest, abdominal, and lower limb trauma should also be investigated for pelvic trauma. Pelvic fractures can be associated with appreciable blood loss, concealed exsanguination, and blood transfusion is often required. In addition, this bleeding tends to form a significant pelvic hematoma, which can compress nerves, press on organs, and inhibit pelvic visceral function, Fig. 625. There are many ways of classifying pelvic fractures, which enable the surgeon to determine the appropriate treatment and the patient's prognosis. Pelvic fractures are generally of 4 types. Type 1 injuries occur without disruption of the bony pelvic ring, e.g., a fracture of the iliac crest. These types of injuries are unlikely to represent significant trauma, though in the case of a fracture of the iliac crest, blood loss needs to be assessed. Type 2 injuries occur with a single break in the bony pelvic ring. An example of this would be a single fracture with diastasis separation of the symphysis pubis. Again, these injuries are relatively benign in nature, but it may be appropriate to assess for blood loss. Continues. In the clinic, Kant had 3 injuries occur with double breaks in the bony pelvic ring. These include bilateral fractures of the pubic rami, which may produce urethral damage, and type 4 injuries occur at and around the acetabulum. Other types of pelvic ring injuries include fractures of the pubic rami and disruption of the sacroiliac joint with or without dislocation. This may involve significant visceral pelvic trauma and hemorrhage. Other general pelvic injuries include stress fractures and insufficiency fractures, as seen in athletes and elderly patients with osteoporosis, respectively. The femur is the bone of the thigh and the longest bone in the body. Its proximal end is characterized by a head and neck, and 2 large projections, the greater and lesser trochanters, on the upper part of the shaft, Figure 626. The head of the femur is spherical and articulates with the acetabulum of the pelvic bone. It is characterized by a non-articular pit fovea on its medial surface for the attachment of the ligament of the head. The neck of the femur is a cylindrical strut of bone that connects the head to the shaft of the femur. It projects supermedially from the shaft at an angle of approximately 125 deg and projects slightly forward. The orientation of the neck relative to the shaft increases the range of movement of the hip joint. The upper part of the shaft of the femur bears a greater and lesser trochanter, which are attachment sites for muscles that move the hip joint. Greater and lesser trochanters. The greater trochanter extends superiorly from the shaft of the femur just lateral to the region where the shaft joins the neck of the femur, Fig. 626. It continues posteriorly where its medial surface is deeply grooved to form the trochanteric fossa. The lateral wall of this fossa bears a proximal femur. Fig. 6.2. 5 multiple fractures of the pelvis. Radiograph with contrast in the bladder. A large accumulation of blood is deforming the bladder. Distinct oval depression for attachment of the obturator externus muscle. The greater trochanter has an elongate ridge on its anterolateral surface for attachment of the gluteus minimus, and a similar ridge more posteriorly on its lateral surface for attachment of the gluteus medius. Between these 2 points, the greater trochanter is palpable. On the medial side of the superior aspect of the greater trochanter and just above the trochanteric fossa is a small impression for attachment of the obturator internus and its associated gemelli muscles. And immediately above and behind this feature is an impression on the margin of the trochanter for attachment of the piriformis muscle. The lesser trochanter is smaller than the greater trochanter and has a blunt conical shape. It projects posteromedially from the shaft of the femur just inferior to the junction with the neck, Figure 6.26. It is the attachment site for the combined tendons of psoas major and iliacus muscles. Extending between the 2 trochanters and separating the shaft from the neck of the femur are the intertrochanteric line and intertrochanteric crest. Intertrochanteric line. The intertrochanteric line is a ridge of bone on the anterior surface of the upper margin of the shaft that proximal end of the femur right. surface of the upper intertrochanteric line. The intertrochanteric line is a ridge of bone on the anterior surface of the upper margin of the shaft that proximal end of the femur right, A. Anterior view, B. Medial view, C. Posterior view, D. Lateral view, descends medially from a tubercle on the anterior surface of the base of the greater trochanter to a position just anterior to the base of the lesser trochanter, figure 6.26. It is continuous with the pectineal line, spiral line, which curves medially under the lesser trochanter and around the shaft of the femur to merge with the medial margin of the linea aspera on the posterior aspect of the femur. Intertrochanteric crest. The intertrochanteric crest is on the posterior surface of the femur and descends medially across the bone from the posterior margin of the greater trochanter to the base of the lesser trochanter, figure 6.26. It is a broad, smooth ridge of bone with a prominent tubercle, the quadrate tubercle, on its upper half, which provides attachment for the quadratus femoris muscle. Shaft of the femur. The shaft of the femur descends from lateral to medial in the coronal plane at an angle of 7 degrees from the vertical axis, figure 6.27. The distal end of the femur is therefore closer to the midline than the upper end of the shaft. The middle third of the shaft of the femur is triangular in shape with smooth lateral and medial margins between anterior, lateral, posterolateral, and medial, posteromedial surfaces. The posterior margin is broad and forms a prominent raised crest, the linea aspera. The linea aspera is a major site of muscle attachment in the thigh. In the proximal third of the femur, the medial and lateral margins of the linea aspera diverge and continue superiorly as the pectineal line and gluteal tuberosity, respectively figure 6.27. And the pectineal line curves anteriorly under the lesser trochanter and joins the intertrochanteric line. The gluteal tuberosity is a broad linear roughening that curves laterally to the base of the greater trochanter. The gluteus maximus muscle is attached to the gluteal tuberosity. The triangular area enclosed by the pectineal line, the gluteal tuberosity, and the intertrochanteric crest is the posterior surface of the proximal end of the femur. In the clinic, femoral neck fractures. Femoral neck fractures, figure 6.666, interrupt the blood supply to the femoral head. The blood supply to the head and neck is primarily from an arterial ring formed by the branches of the medial and lateral circumflex femoral arteries around the base of the femoral neck. From here, vessels course along the neck, penetrate the capsule, and supply the femoral head. The blood supply to the femoral head and femoral neck is further enhanced by the artery of the ligamentum teres, a branch of the obturator artery, which is generally small and variable. Femoral neck fractures may disrupt associated vessels and lead to necrosis of the femoral head. Femoral neck fractures can be divided into 3 categories depending on the location of the fracture line. Subcapital fracture line passes across the femoral head, neck junction. Transcervical fracture line passes through the mid-portion of the femoral neck, and basicervical fracture line passes across the base of the neck. Subcapital fractures have the highest risk of developing necrosis of the femoral head, and basicervical fractures have the lowest risk. Elderly patients with osteoporosis tend to have transverse subcapital fractures following low-energy trauma, such as a fall from a standing height. Conversely, younger patients usually sustain more vertical fractures of the distal femoral neck, basicervical, after high-energy trauma such as a fall from a great height or due to axial load applied to an abducted knee, such as during a motor vehicle accident. Fractured neck of femur, figure 6.28. This radiograph of the pelvis, antero-posterior view, demonstrates a fracture of the neck of the femur. In the clinic, intertrochanteric fractures. In these fractures, the break usually runs from the greater trochanter through to the lesser trochanter and does not involve the femoral neck. Intertrochanteric fractures preserve the femoral neck blood supply and do not render the femoral head ischemic. They are most commonly seen in the elderly and result from low energy impact, Fig. 629. Sometimes isolated fractures of the greater or the lesser trochanter can occur. An isolated fracture of the lesser trochanter in adults is most commonly pathological and due to an underlying malignant deposit. In the clinic, femoral shaft fractures. An appreciable amount of energy is needed to fracture the femoral shaft. This type of injury is therefore accompanied by damage to the surrounding soft tissues, which include the muscle compartments and the structures they contain. Hip joint. The hip joint is a synovial articulation between the head of the femur and the acetabulum of the pelvic bone, figure 6.30a. The joint is a multiaxial ball and socket joint designed for stability and weight bearing at the expense of mobility. Movements at the joint include flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction. When considering the effects of muscle action on the hip joint, the long neck of the femur and the angulation of the neck on the shaft of the femur must be borne. Fig. 6.29. Antero-posterior radiograph showing an intertrochanteric fracture of proximal end of femur. In mind, for example, medial and lateral rotation of the femur involves muscles that move the greater trochanter forward and backward respectively. Relative to the acetabulum, figure 6.30b, the articular surfaces of the hip joint are the spherical head of the femur and the lunate surface of the acetabulum of the pelvic bone. The acetabulum almost entirely encompasses the hemispherical head of the femur and contributes substantially to joint stability. The non-articular acetabular fossa contains loose connective tissue. The lunate surface is covered by hyaline cartilage and is broadest superiorly. Except for the fovea, the head of the femur is also covered by hyaline cartilage. The rim of the acetabulum is raised slightly by a fibrocartilaginous collar, the acetabular labrum. Inferiorly, the labrum bridges across the acetabular notch as the transverse acetabular ligament and converts the notch into a foramen, figure 631a, Fig. 631 hip joint. A. Transverse acetabular ligament. B. Ligament of the head of the femur. The head of the femur has been laterally rotated out of the acetabulum to show the ligament. The ligament of the head of the femur is a flat band of delicate connective tissue that attaches at one end to the fovea on the head of the femur and at the other end to the acetabular fossa, transverse acetabular ligament, and margins of the acetabular notch, Fig. 631b. It carries a small branch of the obturator artery, which contributes to the blood supply of the head of the femur. The synovial membrane attaches to the margins of the articular surfaces of the femur and acetabulum, forms a tubular covering around the ligament of the head of the femur, and lines the fibrous membrane of the joint Figs. 631b and 632. From its attachment to the margin of the head of the femur, the synovial membrane covers the neck of the femur before reflecting onto the fibrous membrane, figure 6.32. The fibrous membrane that encloses the hip joint is strong and generally thick. Medially, it is attached to the margin of the acetabulum, the transverse acetabular ligament, and the adjacent margin of the obturator foramen, Fig. 633a. Laterally, it is attached to the intertrochanteric line on the anterior aspect of the femur and to the neck of the femur just proximal to the intertrochanteric crest on the posterior surface. Fig. 6.3. Fibrous membrane and ligaments of the hip joint. A. Fibrous membrane of the joint capsule, anterior view. B. Iliofemoral and pubofemoral ligaments, anterior view. C. Ischiofemoral ligament, posterior view, ligaments. 3 ligaments reinforce the external surface of the fibrous membrane and stabilize the joint, the iliofemoral, pubofemoral, and ischiofemoral ligaments. The iliofemoral ligament is anterior to the hip joint and is triangular shaped, Fig. 633b. Its apex is attached to the ilium between the anterior inferior iliac spine and the margin of the acetabulum, and its base is attached along the intertrochanteric line of the femur. Parts of the ligament attached above and below the intertrochanteric line are thicker than the part attached to the central part of the line. This results in the ligament having a Y appearance. The pubofemoral ligament is antero-inferior to the hip joint, figure 6.33b. It is also triangular in shape, with its base attached medially to the iliopubic eminence, adjacent bone, and obturator membrane. Laterally, it blends with the fibrous membrane and with the deep surface of the iliofemoral ligament. The ischiofemoral ligament reinforces the posterior aspect of the fibrous membrane, figure 6.333c. It is attached medially to the ischium, just posterior-inferior to the acetabulum, and laterally to the greater trochanter, deep to the iliofemoral ligament. The fibers of all three ligaments are oriented in a spiral fashion around the hip joint so that they become taut when the joint is extended. This stabilizes the joint and reduces the amount of muscle energy required to maintain a standing position. Vascular supply to the hip joint is predominantly through branches of the obturator artery, medial and lateral circumflex femoral arteries, superior and inferior gluteal arteries, and the first perforating branch of the deep artery of the thigh. The articular branches of these vessels form a network around the joint, fig 634. The hip joint is innervated by articular branches from the femoral, obturator, and superior gluteal nerves, and the nerve to the quadratus femoris, gateways to the lower limb. There are four major routes by which structures pass from the abdomen and pelvis into and out of the lower limb. These are the obturator canal, the greater sciatic foramen, the lesser sciatic foramen, and the gap between the inguinal ligament and the anterosuperior margin of the pelvis, fig 635, obturator canal. The obturator canal is an almost vertically oriented passageway at the anterosuperior edge of the obturator foramen, fig. It is bordered above by a groove, obturator groove, on the inferior surface of the superior ramus of the pubic bone, and below by the upper margin of the obturator membrane, which fills most of the obturator foramen, and by muscles obturator internus and externus attached to the inner and outer surfaces of the obturator membrane and surrounding bone. The obturator canal connects the abdominopelvic region with the medial compartment of the thigh. The obturator nerve and vessels pass through the canal. Greater sciatic foramen. The greater sciatic foramen is formed on the posterolateral pelvic wall and is the major route for structures to pass between the pelvis and the gluteal region of the lower limb, fig 630. The margins of the foramen are formed by the greater sciatic notch on parts of the upper borders of the sacrospinous and sacrotuberous ligaments and on the lateral border of the sacrum. The piriformis muscle passes out of the pelvis into the gluteal region through the greater sciatic foramen and separates the foramen into two parts, a part above the muscle and a part below. The superior gluteal nerve and vessels pass through the greater sciatic foramen above the piriformis, when the sciatic nerve, inferior gluteal nerve and vessels, pudendal nerve and internal pudendal vessels, posterior cutaneous nerve of the thigh, nerve to the obturator internus and gemellus superior, and nerve to the quadratus femoris and gemellus inferior pass through the greater sciatic foramen below the muscle, lesser sciatic foramen. The lesser sciatic foramen is inferior to the greater sciatic foramen on the posterolateral pelvic wall, fig 635. It is also inferior to the lateral attachment of the pelvic floor, levator ani and coccygeus muscles to the pelvic wall, and therefore connects the gluteal region with the perineum. A tendon of the obturator internus passes from the lateral pelvic wall through the lesser sciatic foramen into the gluteal region to insert on the femur, the pudendal nerve and internal pudendal vessels, which first exit the pelvis by passing through the greater sciatic foramen below the piriformis muscle, enter the perineum below the pelvic floor, by passing around the ischial spine and sacrospinous ligament, and medially through the lesser sciatic foramen, gap between the inguinal ligament and pelvic bone. The large crescent-shaped gap between the inguinal ligament above and the anterosuperior margin of the pelvic bone below is the major route of communication between the abdomen and the anteromedial aspect of the thigh, figure 6.35. The psoas major, iliacus, and pectineus muscles pass through this gap to insert onto the femur. The major blood vessels, femoral artery and vein, and lymphatics of the lower limb also pass through it, as does the femoral nerve, to enter the femoral triangle of the thigh. Nerves that enter the lower limb from the abdomen and pelvis are terminal branches of the lumbosacral plexus on the posterior wall of the abdomen and the posterior lateral walls of the pelvis, figures 6.36 and table 6.1. The lumbar plexus is formed by the anterior rami of spinal nerves, loaned to L3 and part of L4, see Chapter 4, pp. 398-401. The rest of the anterior ramus of L4 and the anterior ramus of L5 combine to form the lumbosacral trunk, which enters the pelvic cavity and joins with the anterior rami of S1 to S3 and part of S4 to form the sacral plexus. See Chapter 5, pp. 480-486. Major nerves that originate from the lumbosacral plexus and leave the abdomen and pelvis to enter the lower limb include the femoral nerve, obturator nerve, sciatic nerve, superior gluteal nerve, and inferior gluteal nerve. Other nerves that also originate from the plexus and enter the lower limb to supply skin or muscle include the lateral cutaneous nerve of the thigh, nerve to the obturator internus, nerve to the quadratus femoris, posterior cutaneous nerve of the thigh, perforating cutaneous nerve, and branches of the ilioinguinal and genitofemoral nerves. Femoral nerve. The femoral nerve carries contributions from the anterior rami of L2 to L4 and leaves the abdomen by passing through the gap between the inguinal ligament and superior margin of the pelvis to enter the femoral triangle on the anteromedial aspect of the thigh, Fig. 635 and Table 6.1. In the femoral triangle, it is lateral to the femoral artery. The femoral nerve innervates all muscles in the anterior compartment of the thigh. In the abdomen, gives rise to branches that innervate the iliacus and pectineus muscles and innervates skin over the anterior aspect of the thigh, the anteromedial side of the knee, the medial side of the leg, and the medial side of the foot. Table 6.1 branch ilioinguinal genitofemoral femoral obturator branches of the lumbosacral plexus associated with the lower limb spinal segments lone function. Motor no motor function in lower limb but innervates muscles of the abdominal wall. No motor function in lower limb but genital branch. Innervates cremaster muscle in the wall of the spermatic cord. In men, lone L2 to L4. All muscles in the anterior compartment of thigh. In the abdomen, also gives rise to branches that supply iliacus and pectineus L2 to L4. All muscles in the medial compartment of thigh, except pectinus and the part of adductor magnus attached to the ischium. Also innervates obturator externus function. Sensory cutaneous skin over, anteromedial part of upper thigh, and adjacent skin of perineum femoral branch. Innervates skin on anterior central part of upper thigh. The genital branch innervates skin and anterior part of perineum, anterior scrotum in men, in mons pubis and anterior labia majora. In women, skin over the anterior thigh, anteromedial knee, medial side of the leg, and the medial side of the foot, skin over upper medial aspect of thigh. Table 6.1 branches of the lumbosacral plexus associated with the lower limb. Cont branch sciatic superior gluteal, inferior gluteal, lateral cutaneous, nerve of thigh posterior, cutaneous nerve of thigh, nerve to quadratus femoris, nerve to obturator internus, perforating cutaneous nerve spinal segments L4 to S3, L4 to S1 L5 to S2 L2, L3 S1 to S3 L4 to S1 L5 to S2 S2, S3 function motor all muscles in posterior compartment of thigh. and the part of adductor magnus attached to the ischium. All muscles in the leg and foot muscles of the gluteal region, gluteus medius, gluteus minimus, tensor fasciae latae muscle of the gluteal region, gluteus maximus is muscles of gluteal region quadratus, femoris and gemellus inferior muscles of gluteal region, obturator internus and gemellus superior function, sensory cutaneous skin over lateral side of leg and foot, and over the sole and dorsal surface of foot parietal peritoneum and iliac fossa, skin over anterolateral thigh skin over gluteal, fold and upper medial aspect of thigh and adjacent perineum, posterior aspect of thigh and upper posterior leg skin over medial aspect of gluteal fold, obturator nerve. The obturator nerve, like the femoral nerve, originates from L2 to L4. It descends along the posterior abdominal wall, passes through the pelvic cavity, and enters the thigh by passing through the obturator canal, figure 6 and table. The obturator nerve innervates all muscles in the medial compartment of the thigh, except the part of the adductor magnus muscle that originates from the ischium and the pectineus muscle, which are innervated by the sciatic and the femoral nerves, respectively. The obturator externus muscle and skin on the medial side of the upper thigh. Sciatic nerve. The sciatic nerve is the largest nerve of the body and carries contributions from L4 to S3. It leaves the pelvis through the greater sciatic foramen inferior to the piriformis muscle, enters and passes through the gluteal region, Fig 636 and Table 6.1, and then enters the posterior compartment of the thigh where it divides into its two major branches, the common fibular nerve and metibial nerve. Posterior divisions of L4 to S2 are carried in the common fibular part of the nerve, and the anterior divisions of L4 to S3 are carried in the tibial part. The sciatic nerve innervates all muscles in the posterior compartment of the thigh. The part of the adductor magnus originating from the ischium in all muscles in the leg and foot, and skin on the lateral side of the leg and the lateral side and sole of the foot. Gluteal nerves. The gluteal nerves are major motor nerves of the gluteal region. The superior gluteal nerve, Fig 636 and Table 6.1, carries contributions from the anterior rami of L4 to S1, leaves the pelvis through the greater sciatic foramen above the piriformis muscle, and innervates the gluteus medius and minimus muscles, and the tensor fasciae latae muscle. The inferior gluteal nerve, Fig 636 and Table 6.1, is formed by contributions from L5 to S2, leaves the pelvis through the greater sciatic foramen inferior to the piriformis muscle, and enters the gluteal region to supply the gluteus maximus, ilioinguinal, and genitofemoral nerves. Terminal sensory branches of the ilioinguinal nerve L1 and the genitofemoral nerve L1 L2 descend into the upper thigh from the lumbar plexus. The ilioinguinal nerve originates from the superior part of the lumbar plexus, descends around the abdominal wall in the plane between the transversus, abdominis, and internal oblique muscles, and then passes through the inguinal canal to leave the abdominal wall through the superficial inguinal ring, 636 and Table 6.1. Its terminal branches innervate skin on the medial side of the upper thigh and adjacent parts of the perineum. The genitofemoral nerve passes anteroinferiorly through the psoas major muscle on the posterior abdominal wall and descends on the anterior surface of the psoas major, Fig 636 and Table 6.1. Its genital branch innervates anterior aspects of the perineum. Its femoral branch passes into the thigh by crossing under the inguinal ligament, where it is lateral to the femoral artery. It passes superficially to innervate skin over the upper central part of the anterior thigh. Lateral cutaneous nerve of thigh. The lateral cutaneous nerve of the thigh originates from L2 and L3. It leaves the abdomen either by passing through the gap between the inguinal ligament and the pelvic bone just medial to the anterior superior iliac spine, or by passing directly through the inguinal ligament, Fig 636 and Table 6.1, it supplies skin on the lateral side of the thigh. Nerve 2 quadratus femoris and nerve 2 obturator internus. The nerve to the quadratus femoris L4 to S1 and the nerve to the obturator internus L5 to S2 are small motor nerves that originate from the sacral plexus. Both nerves pass through the greater sciatic foramen inferior to the piriformis muscle and enter the gluteal region, Fig 636 and Table 6.1. The nerve to the obturator internus supplies the gemellus superior muscle in the gluteal region and then loops around the ischial spine and enters the perineum through the lesser sciatic foramen to penetrate the perineal surface of the obturator internus muscle. The nerve to the quadratus femoris supplies the gemellus inferior and quadratus femoris muscles, posterior cutaneous nerve of thigh. The posterior cutaneous nerve of the thigh is formed by contributions from S1 to S3 and leaves the pelvic cavity through the greater sciatic foramen inferior to the piriformis muscle, Figure 6.36 and Table 6.1. It passes vertically through the gluteal region deep to the gluteus maximus and enters the posterior thigh and innervates a longitudinal band of skin over the posterior aspect of the thigh that continues into the upper leg and skin over the gluteal fold over the upper medial part of the thigh and the adjacent regions of the perineum. Perforating cutaneous nerve. The perforating cutaneous nerve is a small sensory nerve formed by contributions from S2 and S3. It leaves the pelvic cavity by penetrating directly through the sacrotuberous ligament, Fig 636 and Table 6.1, and passes inferiorly around the lower border of the gluteus maximus, where it overlaps with the posterior cutaneous nerve of the thigh in innervating skin over the medial aspect of the gluteal fold. Arteries. Femoral artery. The major artery supplying the lower limb is the femoral artery, Figure 6.37, which is the continuation of the external iliac artery in the abdomen. The external iliac artery becomes the femoral artery as the vessel passes under the inguinal ligament to enter the femoral triangle in the anterior aspect of the thigh. Branches supply most of the thigh and all of the leg and foot. Superior and inferior gluteal arteries in the obturator artery. Other vessels supplying parts of the lower limb include the superior and inferior gluteal arteries and the obturator artery, Fig 637. The superior and inferior gluteal arteries originate in the pelvic cavity as branches of the internal iliac artery. See Chapter 5, pp. 489 to 492, and supply the gluteal region. The superior gluteal artery leaves the pelvis through the greater sciatic foramen above the piriformis muscle, and the inferior gluteal artery leaves through the same foramen, but below the piriformis muscle. The obturator artery is also a branch of the internal iliac artery in the pelvic cavity. See Chapter 5, pp. 494-91. And passes through the obturator canal to enter and supply the medial compartment of the thigh. Branches of the femoral, inferior gluteal, superior gluteal, and obturator arteries, together with branches from the internal pudendal artery of the perineum, interconnect to form an anastomotic network in the upper thigh and gluteal region. The presence of these anastomotic channels may provide collateral circulation. When one of the vessels is interrupted, veins draining the lower limb form superficial and deep groups. The deep veins generally follow the arteries femoral, superior gluteal, inferior gluteal, and obturator. The major deep vein draining the limb is the femoral vein, Figure 6.38. It becomes the external iliac vein when it passes under the inguinal ligament to enter the abdomen. The superficial veins are in the subcutaneous connective tissue and are interconnected with and ultimately drain into the deep veins. The superficial veins form two major channels, the great saphenous vein and the small saphenous vein. Both veins originate from a dorsal venous arch in the foot. The great saphenous vein originates from the medial side of the dorsal venous arch and then ascends up the medial side of the leg, knee, and thigh to connect with the femoral vein just inferior to the inguinal ligament. The small saphenous vein originates from the lateral side of the dorsal venous arch, ascends up the posterior surface of the leg, and then penetrates deep fascia to join the popliteal vein posterior to the knee. Proximal to the knee, the popliteal vein becomes the femoral vein. In the clinic, varicose veins. The normal flow of blood in the lower limbs is from the skin and subcutaneous tissues to the superficial veins, which drain via perforating veins to the deep veins, which in turn drain into the iliac veins and inferior vena cava. The normal flow of blood in the venous system depends upon the presence of competent valves, which prevent reflux. Venous return is supplemented with contraction of the muscles in the lower limb, which pump the blood toward the heart. When venous valves become incompetent, they tend to place extra pressure on more distal valves, which may also become incompetent. This condition produces dilated, tortuous superficial veins, varicose veins, in the distribution of the great long and small short saphenous venous systems. Varicose veins occur more commonly in women than in men, and symptoms are often aggravated by pregnancy. Some individuals have a genetic predisposition to developing varicose veins. Valves may also be destroyed when a deep vein thrombosis occurs if the clot incorporates the valve into its interstices. During the process of healing and recanalization, the valve is destroyed, rendering it incompetent. Typical sites for valvular incompetence include the junction between the great long saphenous vein and the femoral vein, perforating veins in the mid-thigh, and the junction between the small short saphenous vein and the popliteal vein. Varicose veins may be unsightly, and soft tissue changes may occur with chronic venous incompetence as the venous pressure rises. Increased venular and capillary pressure damages the cells, and blood products extrude into the soft tissue. This may produce a brown pigmentation in the skin, and venous eczema may develop. Furthermore, if the pressure remains high, the skin may break down and ulcerate, and many weeks of hospitalization may be needed for this to heal. Treatments for varicose veins include tying off the valve and stripping, removing the great long and small short saphenous systems, in some cases, valvular reconstruction. In the clinic, deep vein thrombosis. Thrombosis may occur in the deep veins of the lower limb and within the pelvic veins. Its etiology was eloquently described by Virchow, who described the classic triad: venous stasis, injury to the vessel wall, and hypercoagulable states that precipitates thrombosis. In some patients, a deep vein thrombosis, DVT, in the calf veins may propagate into the femoral veins. This clot may break off and pass through the heart to enter the pulmonary circulation, resulting in occlusion of the pulmonary artery, cardiopulmonary arrest, and death. A significant number of patients undergoing surgery are likely to develop a DVT, so most surgical patients are given specific prophylactic treatment to prevent thrombosis. A typical DVT prophylactic regimen includes anticoagulant injections and graduated stockings to prevent deep venous stasis and facilitate emptying of the deep veins. Although physicians aim to prevent the formation of DVT, it is not always possible to detect it because there may be no clinical signs. Calf muscle tenderness, postoperative pyrexia, and limb swelling can be helpful clues. The diagnosis is predominantly made by duplex Doppler sonography, or rarely by ascending venography. If DVT is confirmed, intravenous and oral anticoagulation are started to prevent extension of the thrombus. Lymphatics. Most lymphatic vessels in the lower limb drain into superficial and deep inguinal nodes located in the fascia, just inferior to the inguinal ligament. Figure 6639, superficial inguinal nodes. The superficial inguinal nodes, approximately 10 in number, are in the superficial fascia and parallel the course of the inguinal ligament in the upper thigh. Medially, they extend inferiorly along the terminal part of the great saphenous vein. Superficial inguinal nodes receive lymph from the gluteal region, lower abdominal wall, perineum, and superficial regions of the lower limb. They drain via vessels that accompany the femoral vessels into external iliac nodes associated with the external iliac artery in the abdomen. Deep inguinal nodes. The deep inguinal nodes, up to 3 in number, are medial to the femoral vein, figure 6.39. The deep inguinal nodes receive lymph from deep lymphatics associated with the femoral vessels and from the glands penis or clitoris in the perineum. They interconnect with the superficial inguinal nodes and drain to the external iliac nodes via vessels that pass along the medial side of the femoral vein as it passes under the inguinal ligament. The space through which the lymphatic vessels pass under the inguinal ligament is the femoral canal. Popliteal nodes. In addition to the inguinal nodes, there is a small collection of deep nodes posterior to the knee close to the popliteal vessels. Figure 6.39. These popliteal nodes receive lymph from superficial vessels, which accompany the small saphenous vein, and from deep areas of the leg and foot. They ultimately drain into the deep and superficial inguinal nodes, deep fascia, and the saphenous opening, fascia lata. The outer layer of deep fascia in the lower limb forms a thick, stocking-like membrane which covers the limb and lies beneath the superficial fascia, figure 6.40a. This deep fascia is particularly thick in the thigh and gluteal region and is termed the fascia lata. The fascia lata is anchored superiorly to bone and soft tissues along a line of attachment that defines the upper margin of the lower limb. Beginning anteriorly and circling laterally around the limb, this line of attachment includes the inguinal ligament, iliac crest, sacrum coccyx, sacrotuberous ligament, inferior ramus of the pubic bone, body of the pubic bone, and superior ramus of the pubic bone. Inferiorly, the fascia lata is continuous with the deep fascia of the leg, iliotibial tract. The fascia lata is thickened laterally into a longitudinal band, the iliotibial tract, which descends along the lateral margin of the limb from the tuberculum of the iliac crest to a bony attachment just below the knee, figure 6.40b. The superior aspect of the fascia lata in the gluteal region splits anteriorly to enclose the tensor fasciae latae muscle and posteriorly to enclose the gluteus maximus muscle. One in the tensor fasciae latae muscle is partially enclosed by and inserts into the superior and anterior aspects of the iliotibial tract. Figure 6.40 fascia lata. A. Right limb, anterior view. B. Lateral view. Most of the gluteus maximus muscle inserts into the posterior aspect of the iliotibial tract. The tensor fasciae latae and gluteus maximus muscles, working through their attachments to the iliotibial tract, hold the leg in extension once other muscles have extended the leg at the knee joint. The iliotibial tract and its two associated muscles also stabilize the hip joint by preventing lateral displacement of the proximal end of the femur away from the acetabulum, saphenous opening. The fascia lata has one prominent aperture on the anterior aspect of the thigh just inferior to the medial end of the inguinal ligament, the saphenous opening, which allows the great saphenous vein to pass from superficial fascia through the deep fascia to connect with the femoral vein, figure 6.4. The margin of the saphenous opening is formed by the free medial edge of the fascia lata as it descends from the inguinal ligament and spirals around the lateral side of the great saphenous vein immediately under the femoral vein to attach to the pectineal line, pecten pubis of the pelvic bone. Femoral triangle. The femoral triangle is a wedge-shaped depression formed by muscles in the upper thigh at the junction between the anterior abdominal wall and the lower limb. Figure 6.42. The base of the triangle is the inguinal ligament. The medial border is the medial margin of the adductor longus muscle in the medial compartment of the thigh. The lateral margin is the medial margin of the sartorius muscle in the anterior compartment of the thigh. And the floor of the triangle is formed medially by the pectineus and adductor longus muscles in the medial compartment of the thigh, and laterally by the iliopsoas muscle descending from the abdomen. The apex of the femoral triangle points inferiorly and is continuous with the fascial canal, adductor canal, which descends medially down the thigh and posteriorly through an aperture in the lower end of one of the largest of the adductor muscles in the thigh, the adductor magnus muscle, to open into the popliteal fossa behind the knee. The femoral nerve, artery, and vein and lymphatics pass between the abdomen and lower limb under the inguinal ligament, and in the femoral triangle, figure 6.43, the femoral artery and vein pass inferiorly through the adductor canal and become the popliteal vessels behind the knee, where they meet and are distributed with branches of the sciatic nerve, which descends through the posterior thigh from the gluteal region. From lateral to medial, major structures in the femoral triangle are the femoral nerve, the femoral artery, the femoral vein, and lymphatic vessels. The femoral artery can be palpated in the femoral triangle just inferior to the inguinal ligament and midway between the anterior superior iliac spine and the pubic symphysis. Femoral sheath. In the femoral triangle, the femoral artery and vein and the associated lymphatic vessels are surrounded by a funnel-shaped sleeve of fascia, the femoral sheath. The sheath is continuous superiorly with the transversalis fascia and iliac fascia of the abdomen and merges inferiorly with connective tissue associated with the vessels. Each of the three structures surrounded by the sheath is contained within a separate fascial compartment within the sheath. The most medial compartment, the femoral canal, contains the lymphatic vessels and is conical in shape. The opening of this canal superiorly is potentially a weak point in the lower abdomen and is the site for femoral hernias. The femoral nerve is lateral to and not contained within the femoral sheath in the clinic. Vascular access to the lower limb. Deep and inferior to the inguinal ligament are the femoral artery and femoral vein. The femoral artery is palpable as it passes over the femoral head and may be easily demonstrated using ultrasound. If arterial or venous access is needed rapidly, a physician can use the femoral approach to these vessels. Many radiological procedures involve catheterization of the femoral artery or the femoral vein to obtain access to the contralateral lower limb, the ipsilateral lower limb, the vessels of the thorax and abdomen, and the cerebral vessels. Cardiologists also use the femoral artery to place catheters and vessels around the arch of the aorta and into the coronary arteries to perform coronary angiography and angioplasty. Access to the femoral vein permits catheters to be maneuvered into the renal veins, the gonadal veins, the right atrium, and the right side of the heart, including the pulmonary artery and distal vessels of the pulmonary tree. Access to the superior vena cava and the great veins of the neck is also possible. Fig. 6.43 Contents of the femoral triangle. Gluteal region. The gluteal region lies posterolateral to the bony pelvis and proximal end of the femur. Figure 6.44. Muscles in the region mainly abduct, extend, and laterally rotate the femur relative to the pelvic bone. The gluteal region communicates anteromedially with the pelvic cavity and perineum through the greater sciatic, foramen and lesser sciatic foramen, respectively. Inferiorly, it is continuous with the posterior thigh. The sciatic nerve enters the lower limb from the pelvic cavity by passing through the greater sciatic foramen and descending through the gluteal region into the posterior thigh and then into the leg and foot. Pudendal nerve and internal pudendal vessels pass between the pelvic cavity and perineum by passing first through the greater sciatic foramen to enter the gluteal region and then immediately passing through the lesser sciatic foramen to enter the perineum. The nerve to the obturator internus and gemellus superior follows a similar course. Other nerves and vessels that pass through the greater sciatic foramen from the pelvic cavity supply structures in the gluteal region itself. Muscles. Muscles of the gluteal region, table 6.2, are composed mainly of two groups. A deep group of small muscles, which are mainly lateral rotators of the femur at the hip joint, and include the piriformis, obturator internus, gemellus superior, gemellus inferior, and quadratus femoris, a more superficial group of larger muscles which mainly abduct and extend the hip and include the gluteus minimus, gluteus medius, and gluteus maximus. An additional muscle in this group, the tensor fasciae latae, stabilizes the knee in extension by acting on a specialized longitudinal band of deep fascia, the iliotibial tract, that passes down the lateral side of the thigh to attach to the proximal end of the tibia in the leg. Many of the important nerves in the gluteal region are in the plane between the superficial and deep groups of muscles. Table 6.2, Muscles of the gluteal region. Spinal segments in bold are the major segments innervating the muscle. Muscle piriformis obturator internus gemellus, superior gemellus, inferior quadratus femoris, gluteus minimus, gluteus medius, gluteus maximus, tensor fasciae latae origin, anterior surface of sacrum between anterior sacroforamina, anterolateral wall of true pelvis, deep surface of obturator membrane and surrounding, bone external surface of ischial spine, upper aspect of ischial tuberosity, lateral aspect of the ischium, just anterior to the ischial, tuberosity, external surface of ilium between inferior and anterior gluteal lines, external surface of ilium between anterior and posterior gluteal lines, fascia covering gluteus medius, external surface of ilium behind posterior gluteal line, fascia of erector spinae, dorsal surface of lower sacrum, lateral margin of coccyx, external surface of sacrotuberous ligament, lateral aspect of crest of ilium between, anterior superior iliac spine and tubercle of the crest insertion medial side of superior border of greater trochanter of femur medial, side of greater trochanter of femur, along length of superior surface of the obturator internus tendon and into the medial side of greater trochanter of femur, with obturator internus tendon along length of inferior surface of the obturator internus tendon and into the medial side of greater trochanter of femur, with obturator internus tendon, quadrate tubercle on the intertrochanteric crest of the proximal, femur linear facet on the anterolateral aspect of the greater trochanter, elongate facet on the lateral surface of the greater trochanter, posterior aspect of iliotibial tract of fascia lata, and gluteal tuberosity of proximal femur iliotibial tract of fascia lata innervation branches, from S1 and S2 nerve to obturator internus L5, S1 nerve to obturator internus L5, S1 nerve to quadratus femoris L5, S1 nerve to quadratus femoris L5, S1 superior gluteal nerve L4, L5, S1 superior, gluteal nerve L4, L5, S1, inferior gluteal nerve L5, S1, S2, superior gluteal nerve L4, L5, S1 function, laterally rotates the extended femur at hip joint, abducts flex femur at hip joint, laterally rotates the extended femur at hip joint, abducts flex femur at hip joint, laterally rotates the extended femur at hip joint, abducts flex femur at hip joint, laterally rotates the extended femur at hip joint, abducts flex femur at hip joint, laterally rotates femur at hip joint, abducts femur at hip joint, holds pelvis secure over stance leg and prevents pelvic drop on the opposite swing side during walking, medially rotates thigh, abducts femur at hip joint, holds pelvis secure over stance leg and prevents pelvic drop on the opposite swing side during walking, medially rotates thigh, powerful extensor of flexed femur at hip joint, lateral stabilizer of hip joint and knee joint, laterally rotates and abducts thigh, stabilizes the knee in extension. Deep group, piriformis. The piriformis muscle is the most superior of the deep group of muscles, Fig. 645, and is a muscle of the pelvic wall and of the gluteal region, see Chapter 5, P44. It originates from between the anterior sacral foramina on the anterolateral surface of the sacrum and passes laterally and inferiorly through the greater sciatic foramen. In the gluteal region, the piriformis passes posterior to the hip joint and attaches to a facet on the upper margin of the greater trochanter of the femur. The piriformis externally rotates and abducts the femur at the hip joint and is innervated in the pelvic cavity by the nerve to the piriformis, which originates as branches from S1 and S2 of the sacral plexus See Chapter 5p 485. In addition to its action on the hip joint, the piriformis is an important landmark because it divides the greater sciatic foramen into two regions, one above and one below the piriformis. Vessels and nerves pass between the pelvis and gluteal region by passing through the greater sciatic foramen either above or below the piriformis. Obturator internus. The obturator internus muscle, like the piriformis muscle, is a muscle of the pelvic wall and of the gluteal region, Fig. 645. It is a flat, fan-shaped muscle originating from the medial surface of the obturator membrane, an adjacent bone of the obturator foramen. See Chapter 5 pp 442-443. Because the pelvic floor attaches to a thickened band of fascia across the medial surface of the obturator internus, the obturator internus forms interlateral wall of the pelvic cavity above the pelvic floor and the lateral wall of the ischial fossa in the perineum below the pelvic floor. The muscle fibers of the obturator internus converge to form a tendon, which bends 90 degrees around the ischium between the ischial spine and ischial tuberosity and passes through the lesser sciatic foramen to enter the gluteal region. The tendon then passes postero-inferiorly to the hip joint and attaches to the medial surface of the superior. 568 Figure 6.4. 5 deep muscles in the gluteal region. A. Posterior view. B. Function. Margin of the greater trochanter of the femur just inferior to the attachment of the piriformis muscle. The obturator internus laterally rotates and abducts the femur at the hip joint and is innervated by the nerve to the obturator internus, gemellus superior and inferior. The gemellus superior and inferior, gemelli is Latin for twins, are a pair of triangular muscles associated with the upper and lower margins of the obturator internus tendon, Figure 6.45. The base of the gemellus superior originates from the gluteal surface of the ischial spine. The base of the gemellus inferior originates from the upper gluteal and pelvic surfaces of the ischial tuberosity. Fibers of the gemellus muscles attach along the length of the obturator internus tendon, and the apices of the two muscles insert with the tendon of the obturator internus on the greater trochanter of the femur. The gemellus superior is innervated by the nerve to the obturator internus, and the gemellus inferior is innervated by the nerve to the quadratus femoris. The gemellus muscles act with the obturator internus muscle to laterally rotate and abduct the femur at the hip joint. Quadratus femoris. The quadratus femoris muscle is the most inferior of the deep group of muscles in the gluteal region. Fig. 6. It is a flat, rectangular muscle below the obturator internus muscle and its associated gemellus muscles. The quadratus femoris is attached at one end to a linear roughening on the lateral aspect of the ischium just anterior to the ischial tuberosity and at the other end to the quadrate tubercle on the intertrochanteric crest of the proximal femur. The quadratus femoris laterally rotates the femur at the hip joint and is innervated by the nerve to the quadratus femoris. Superficial group: gluteus minimus and medius. The gluteus minimus and medius muscles are two muscles of the more superficial group in the gluteal region, Figure 6.45. The gluteus minimus is a fan-shaped muscle that originates from the external surface of the expanded upper part of the ilium, between the inferior gluteal line and the anterior gluteal line. The muscle fibers converge inferiorly and laterally to form a tendon, which inserts into a broad linear facet on the anterolateral aspect of the greater trochanter. The gluteus medius overlies the gluteus minimus and is also fan-shaped. It has a broad origin from the external surface of the ilium between the anterior gluteal line and posterior gluteal line, and inserts on an elongate facet on the lateral surface of the greater trochanter. The gluteus medius and minimus muscles abduct the lower limb at the hip joint and reduce pelvic drop over the opposite swing limb during walking by securing the position of the pelvis on the stance limb, Figure 6.45b. Both muscles are innervated by the superior gluteal nerve in the clinic. Trendelenburg's sign. Trendelenburg's sign occurs in people with weak or paralyzed abductor muscles, gluteus medius and gluteus minimus of the hip. The sign is demonstrated by asking the patient to stand on one limb. When the patient stands on the affected limb, the pelvis severely drops over the swing limb. Positive signs are typically found in patients with damage to the superior gluteal nerve. Damage to this nerve may occur with associated pelvic fractures, with space-occupying lesions within the pelvis extending into the greater sciatic foramen, and in some cases, relating to hip surgery during which there has been disruption of and subsequent atrophy of the insertion of the gluteus medius and gluteus minimus tendons on the greater trochanter. In patients with the positive Trendelenburg sign, gait also is abnormal. Typically, during the stance phase of the affected limb, the weakened abductor muscles allow the pelvis to tilt inferiorly over the swing limb. The patient compensates for the pelvic drop by lurching the trunk to the affected side to maintain the level of the pelvis throughout the gait cycle. Gluteus maximus. The gluteus maximus is the largest muscle in the gluteal region and overlies most of the other gluteal muscles, Fig 646. The gluteus maximus is quadrangular in shape and has a broad origin extending from a roughened area of the ilium behind the posterior gluteal line and along the dorsal surface of the lower sacrum and the lateral surface of the coccyx to the external surface of the sacrotuberous ligament. It is also attached to fascia overlying the gluteus medius muscle and, between the ilium and sacrum, to fascia covering the erector spinae muscle, and is often described as being enclosed within 2 layers of the fascia lata, which covers the thigh and gluteal region. Laterally, the upper and superficial lower parts of the gluteus maximus insert into the posterior aspect of a tendinous thickening of the fascia lata, the iliotibial tract, which passes over the lateral surface of the greater trochanter and descends down the thigh and into the upper leg. Deep distal parts of the muscle attached to the elongate gluteal tuberosity of the proximal femur. The gluteus maximus mainly extends the flexed thigh at the hip joint through its insertion into the iliotibial tract. It also stabilizes the knee and hip joints. It is innervated by the inferior gluteal nerve. Tensor fasciae latae. The tensor fasciae latae muscle is the most anterior of the superficial group of muscles in the gluteal region and overlies the gluteus minimus and the anterior part of the gluteus medius, Fig 647. The tensor fasciae latae originates from the outer margin of the iliac crest from the anterior superior iliac spine to approximately the tuberculum of the iliac crest, the muscle. Figure 6.47, tensor fasciae latae. Left gluteal region, lateral view. Fibers descend to insert into the anterior aspect of the iliotibial tract of deep fascia, which runs down the lateral side of the thigh and attaches to the upper tibia. Like the gluteus maximus muscle, the tensor fasciae latae is enclosed within a compartment of the fascia lata. The tensor fasciae latae stabilizes the knee in extension and, working with the gluteus maximus muscle on the iliotibial tract lateral to the greater trochanter, stabilizes the hip joint by holding the head of the femur in the acetabulum, Figure 647. It is innervated by the superior gluteal nerves. 7 nerves enter the gluteal region from the pelvis through the greater sciatic foramen, Figure 6.48. The superior gluteal nerve, sciatic nerve. Nerve to the quadratus femoris. Nerve to the obturator internus. Posterior cutaneous nerve of the thigh, pudendal nerve, and inferior gluteal nerve. An additional nerve, the perforating cutaneous nerve, enters the gluteal region by passing directly through the sacrotuberous ligament. Some of these nerves, such as the sciatic and pudendal nerves, pass through the gluteal region en route to other areas. Nerves such as the superior and inferior gluteal nerves innervate structures in the gluteal region. Many of the nerves in the gluteal region are in the plane between the superficial and deep groups of muscles, superior gluteal nerve. Of all the nerves that pass through the greater sciatic foramen, the superior gluteal nerve is the only one that passes above the piriformis muscle Fig 648. After entering the gluteal region, the nerve loops up over the inferior margin of the gluteus minimus and travels anteriorly and laterally in the plane between the gluteus minimus and medius muscles. The superior gluteal nerve supplies branches to the gluteus minimus and medius muscles and terminates by innervating the tensor fascia latae muscle. Sciatic nerve. The sciatic nerve enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle, figure 6.48. It descends in the plane between the superficial and deep group of gluteal region muscles, crossing the posterior surfaces of first the obturator internus and associated gemellus muscles and then the quadratus femoris muscle. It lies just deep to the gluteus maximus at the midpoint between the ischial tuberosity and the greater trochanter. At the lower margin of the quadratus femoris muscle, the sciatic nerve enters the posterior thigh. The sciatic nerve is the largest nerve in the body and innervates all muscles in the posterior compartment of the thigh that flex the knee and all muscles that work the ankle and foot. It also innervates a large area of skin in the lower limb. Nerve to quadratus femoris. The nerve to the quadratus femoris enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle and deep to the sciatic nerve, Fig 648. Unlike other nerves in the gluteal region, the nerve to the quadratus femoris lies anterior to the plane of the deep muscles. The nerve to the quadratus femoris descends along the ischium deep to the tendon of the obturator internus muscle and associated gemellus muscles to penetrate and innervate the quadratus femoris. It supplies a small branch to the gemellus inferior. Nerve to obturator internus. The nerve to the obturator internus enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle and between the posterior cutaneous nerve of the thigh and the pudendal nerve, Fig 648. It supplies a small branch to the gemellus superior and then passes over the ischial spine and through the lesser sciatic foramen to innervate the obturator internus muscle from the medial surface of the muscle in the perineum. Posterior cutaneous nerve of the thigh. The posterior cutaneous nerve of the thigh enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle and immediately medial to the sciatic nerve, Fig 648. It descends through the gluteal region just deep to the gluteus maximus and enters the posterior thigh. The posterior cutaneous nerve of the thigh has a number of gluteal branches, which loop around the lower margin of the gluteus maximus muscle to innervate skin over the gluteal fold. A small perineal branch passes medially to contribute to the innervation of the skin of the scrotum, or labia majora, in the perineum. The main trunk of the posterior cutaneous nerve of the thigh passes inferiorly, giving rise to branches that innervate the skin on the posterior thigh and leg. Pudendal nerve. The pudendal nerve enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle and medial to the sciatic nerve, figure 6.48. It passes over the sacrospinous ligament and immediately passes through the lesser sciatic foramen to enter the perineum. The course of the pudendal nerve in the gluteal region is short, and the nerve is often hidden by the overlying upper margin of the sacrotuberous ligament. The pudendal nerve is the major somatic nerve of the perineum and has no branches in the gluteal region. Inferior gluteal nerve. The inferior gluteal nerve enters the gluteal region through the greater sciatic foramen inferior to the piriformis muscle and along the posterior surface of the sciatic nerve, figure 6.48. It penetrates and supplies the gluteus maximus muscle, perforating cutaneous nerve. The perforating cutaneous nerve is the only nerve in the gluteal region that does not enter the area through the greater sciatic foramen. It is a small nerve that leaves the sacral plexus in the pelvic cavity by piercing the sacrotuberous ligament. It then loops around the lower border of the gluteus maximus to supply the skin over the medial aspect of the gluteus maximus, Fig 648. In the clinic, Intramuscular injections. From time to time, it is necessary to administer drugs intramuscularly, that is, by direct injection into muscles. This procedure must be carried out without injuring neurovascular structures. A typical site for an intramuscular injection is the gluteal region. The sciatic nerve passes through this region and needs to be avoided. The safest place to inject is the upper outer quadrant of either gluteal region. The gluteal region can be divided into quadrants by two imaginary lines positioned using palpable bony landmarks. Figure 6.49. One line descends vertically from the highest point of the iliac crest. Another line is horizontal and passes through the first line midway between the highest point of the iliac crest and the horizontal plane through the ischial tuberosity. It is important to remember that the gluteal region extends as far forward as the anterior superior iliac spine. The sciatic nerve curves through the upper lateral corner of the lower medial quadrant and descends along the medial margin of the lower lateral quadrant. Occasionally, the sciatic nerve bifurcates into its tibial and common fibular branches in the pelvis, in which case the common fibular nerve passes into the gluteal region through or even above the piriformis muscle. The superior gluteal nerve and vessels normally enter the gluteal region above the piriformis and pass superiorly and forward. The anterior corner of the upper lateral quadrant is normally used for injections to avoid injuring any part of the sciatic nerve or other nerves and vessels in the gluteal region. A needle placed in this region enters the gluteus medius anterosuperior to the margin of the gluteus maximus. Fig. 649 site for intramuscular injections in the gluteal region. Arteries. Two arteries enter the gluteal region from the pelvic cavity through the greater sciatic foramen, the inferior gluteal artery, and the superior gluteal artery. Figure 6.5 are they supply structures in the gluteal region and posterior thigh and have important collateral anastomosis with branches of the femoral artery. Inferior gluteal artery. The inferior gluteal artery originates from the anterior trunk of the internal iliac artery in the pelvic cavity. It leaves the pelvic cavity with the inferior gluteal nerve through the greater sciatic foramen inferior to the piriformis muscle. Fig. 650. The inferior gluteal artery supplies adjacent muscles and descends through the gluteal region and into the posterior thigh, where it supplies adjacent structures and anastomosis with perforating branches of the femoral artery. It also supplies a branch to the sciatic nerve. Superior gluteal artery. The superior gluteal artery originates from the posterior trunk of the internal iliac artery in the pelvic cavity. It leaves the pelvic cavity with the superior gluteal nerve through the greater sciatic foramen above the piriformis muscle. Fig. 650. In the gluteal region, it divides into a superficial branch and a deep branch. The superficial branch passes onto the deep surface of the gluteus maximus muscle. The deep branch passes between the gluteus medius and minimus muscles. In addition to adjacent muscles, the superior gluteal artery contributes to the supply of the hip joint. Branches of the artery also anastomose with the lateral and medial femoral circumflex arteries from the deep femoral artery in the thigh and with the inferior gluteal artery. Figure 6.51. Fig. 6.51 Anastomoses between gluteal arteries and vessels originating from the femoral artery in the thigh. Posterior view. Fig. 6.5 Arteries of the gluteal region. Veins. Inferior and superior gluteal veins follow the inferior and superior gluteal arteries into the pelvis, where they join the pelvic plexus of veins. Peripherally, the veins anastomose with superficial gluteal veins, which ultimately drain anteriorly into the femoral vein. Lymphatics, deep lymphatic vessels of the gluteal region, accompany the blood vessels into the pelvic cavity and connect with internal iliac nodes. Superficial lymphatics drain into the superficial inguinal nodes on the anterior aspect of the thigh. Thigh. The thigh is the region of the lower limb that is approximately between the hip and knee joints. Fig. 652. Anteriorly, it is separated from the abdominal wall by the inguinal ligament. and posteriorly it is separated from the gluteal region by the gluteal fold superficially, and by the inferior margins of the gluteus maximus and quadratus femoris on deeper planes. Structures enter and leave the top of the thigh by 3 roots. Posteriorly, the thigh is continuous with the gluteal region, and the major structure passing between the 2 regions is the sciatic nerve. Anteriorly, the thigh communicates with the abdominal cavity through the aperture between the inguinal ligament and pelvic bone and major structures. Passing through this aperture are the iliopsoas and pectineus muscles, the femoral nerve, artery, and vein and lymphatic vessels. Figure 6.52 thigh. A. Posterior view. B. Anterior view. C. Cross-section through the mid-thigh. In medially, structures including the obturator nerve and associated vessels pass between the thigh and pelvic cavity through the obturator canal. Lower limb. The thigh is divided into 3 compartments by intermuscular septa between the posterior aspect of the femur and the fascia lata, the thick layer of deep fascia that completely surrounds or invests the thigh. Figure 6.52c. The anterior compartment of the thigh contains muscles that mainly extend the leg at the knee joint. The posterior compartment of the thigh contains muscles that mainly extend the thigh at the hip joint and flex the leg at the knee joint. The medial compartment of the thigh consists of muscles that mainly adduct the thigh at the hip joint. The sciatic nerve innervates muscles in the posterior compartment of the thigh. The femoral nerve innervates muscles in the anterior compartment of the thigh, and the obturator nerve innervates most muscles in the medial compartment of the thigh. The major artery, vein, and lymphatic channels enter the thigh anterior to the pelvic bone and pass through the femoral triangle inferior to the inguinal ligament. Vessels and nerves passing between the thigh and leg pass through the popliteal fossa posterior to the knee joint. Bones. The skeletal support for the thigh is the femur. Most of the large muscles in the thigh insert into the proximal ends of the 2 bones of the leg, tibia and fibula, and flex and extend the leg at the knee joint. The distal end of the femur provides origin for the gastrocnemius muscles, which are predominantly in the posterior compartment of the leg and plantarflex the foot. Shaft and distal end of femur. The shaft of the femur is bowed forward and has an oblique course from the neck of the femur to the distal end. Fig. As a consequence of this oblique orientation, the knee is close to the midline under the body's center of gravity. The middle part of the shaft of the femur is triangular in cross-section, figure 6.6-5.3d. In the middle part of the shaft, the femur has smooth medial posteromedial, lateral posterolateral, and anterior surfaces and medial, lateral, and posterior borders. The medial and lateral borders are rounded, whereas the posterior border forms a broad roughened crest, the linea aspera. In proximal and distal regions of the femur, the linea aspera widens to form an additional posterior surface. At the distal end of the femur, this posterior surface forms the floor of the popliteal fossa, and its margins form the medial and lateral supracondylar lines. The medial supracondylar line terminates at a prominent tubercle, the adductor tubercle, on the superior aspect of the medial condyle, a distal end. Just lateral to the lower end of the medial supracondylar line is an elongate roughened area of bone for the proximal attachment of the medial head of the gastrocnemius muscle, figure 6.52. The distal end of the femur is characterized by 2 large condyles, which articulate with the proximal head of the tibia. The condyles are separated posteriorly by an intercondylar fossa and are joined interiorly where they articulate with the patella. The surfaces of the condyles that articulate with the tibia are rounded posteriorly and become flatter inferiorly. On each condyle, a shallow oblique groove separates the surface that articulates with the tibia from the more anterior surface that articulates with the patella. The surfaces of the medial and lateral condyles that articulate with the patella form a V-shaped trench which faces anteriorly. The lateral surface of the trench is larger and steeper than the medial surface. The walls of the intercondylar fossa bear two facets for the superior attachment of the cruciate ligaments, which stabilize the knee joint, figure 653. The wall formed by the lateral surface of the medial condyle has a large oval facet, which covers most of the inferior half of the wall, for attachment of the proximal end of the posterior cruciate ligament. The wall formed by the medial surface of the lateral condyle has a posterior-superior smaller oval facet for attachment of the proximal end of the anterior cruciate ligament. Epicondyles for the attachment of collateral ligaments of the knee joint are bony elevations on the non-articular outer surfaces of the condyles, Fig. 653. Two facets separated by a groove are just posterior to the lateral epicondyle. The upper facet is for attachment of the lateral head of the gastrocnemius muscle. The inferior facet is for attachment of the popliteus muscle. The tendon of the popliteus muscle lies in the groove separating the two facets. The medial epicondyle is a rounded eminence on the medial surface of the medial condyle. Just posterior-superior to the medial epicondyle is the adductor tubercle. Patella. The patella kneecap is the largest sesamoid bone, a bone formed within the tendon of a muscle in the body, and is formed within the tendon of the quadriceps femoris muscle as it crosses anterior to the knee joint to insert on the tibia. The patella is triangular. Its apex is pointed inferiorly for attachment to the patellar ligament, which connects the patella to the tibia, Fig. 654. Its base is broad and thick for the attachment of the quadriceps tendon from above. Its posterior surface articulates with the femur and has medial and lateral facets, which slope away from a raised smooth ridge. The lateral facet is larger than the medial facet for articulation, with the larger corresponding surface on the lateral condyle of the femur. Fig. 654 patella. A. Anterior view. B. Posterior view. C. Superior view. Proximal end of tibia. The tibia is the medial and larger of the two bones in the leg, and is the only one that articulates with the femur at the knee joint. The proximal end of the tibia is expanded in the transverse plane for weight bearing and consists of a medial condyle and a lateral condyle, which are both flattened in the horizontal plane and overhang the shaft, figure 6.55. The superior surfaces of the medial and lateral condyles are articular and separated by an intercondylar region, which contains sites of attachment for strong ligaments, cruciate ligaments, and interarticular cartilages, menisci of the knee joint. The articular surfaces of the medial and lateral condyles and the intercondylar region together form a tibial plateau, which articulates with and is anchored to the distal end of the femur. Inferior to the condyles on the proximal part of the shaft is a large tibial tuberosity and roughenings for muscle and ligament attachments, tibial condyles, and intercondylar areas. The tibial condyles are thick horizontal discs of bone attached to the top of the tibial shaft, Fig. 655. The medial condyle is larger than the lateral condyle and is better supported over the shaft of the tibia. Its superior surface is oval for articulation with the medial condyle. Fig. 6.55, proximal end of the tibia. A. Superior view, tibial plateau. B. Anterior view. C. Posterior view. D. Cross-section through the shaft of tibia of the femur. The articular surface extends laterally onto the side of the raised medial intercondylar tubercle. The superior surface of the lateral condyle is circular and articulates above with the lateral condyle of the femur. The medial edge of this surface extends onto the side of the lateral intercondylar tubercle. The superior articular surfaces of both the lateral and medial condyles are concave, particularly centrally. The outer margins of the surfaces are flatter and are the regions in contact with the interarticular discs, menisci of fibrocartilage in the knee joint. The non-articular posterior surface of the medial condyle bears a distinct horizontal groove for part of the attachment of the semimembranosus muscle, and the undersurface of the lateral condyle bears a distinct circular facet for articulation with the proximal head of the fibula. The intercondylar region of the tibial plateau lies between the articular surfaces of the medial and lateral condyles, figure 6.55. It is narrow centrally, where it is raised to form the intercondylar eminence, sides of which are elevated further to form medial and lateral intercondylar tubercles. The intercondylar region bears 6 distinct facets for the attachment of menisci and cruciate ligaments. The anterior intercondylar area widens anteriorly and bears 3 facets. The most anterior facet is for attachment of the anterior end horn of the medial meniscus. Immediately posterior to the most anterior facet is a facet for the attachment of the anterior cruciate ligament. A small facet for the attachment of the anterior end horn of the lateral meniscus is just lateral to the site of attachment of the anterior cruciate ligament. The posterior intercondylar area also bears 3 attachment facets. The most anterior is for attachment of the posterior horn of the lateral meniscus. Posteromedial to the most anterior facet is the site of attachment for the posterior horn of the medial meniscus. Behind the site of attachment for the posterior horn of the medial meniscus is a large facet for the attachment of the posterior cruciate ligament. In addition to these 6 sites of attachment for menisci and cruciate ligaments, a large anterolateral region of the anterior intercondylar area is roughened and perforated by numerous small nutrient foramina for blood vessels. This region is continuous with a similar surface on the front of the tibia above the tuberosity and lies against infrapatellar connective tissue. Tibial tuberosity. The tibial tuberosity is a palpable inverted triangular area on the anterior aspect of the tibia below the site of junction between the 2 condyles, figure 6.55. It is the site of attachment for the patellar ligament, which is a continuation of the quadriceps femoris tendon below the patella, shaft of tibia. The shaft of the tibia is triangular in cross-section and has 3 surfaces, posterior, medial, and lateral, and 3 borders, anterior, interosseous, and medial, figure 6.55d. The anterior border is sharp and descends from the tibial tuberosity where it is continuous superiorly with a ridge that passes along the lateral margin of the tuberosity and onto the lateral condyle. 1. The interosseous border is a subtle vertical ridge that descends along the lateral aspect of the tibia from the region of bone anterior and inferior to the articular facet for the head of the fibula. The medial border is indistinct superiorly, where it begins at the anterior end of the groove on the posterior surface of the medial tibial condyle, but is sharp in midshaft. The large medial surface of the shaft of the tibia, between the anterior and medial borders, is smooth and subcutaneous and is palpable along almost its entire extent. Medial and somewhat inferior to the tibial tuberosity, this medial surface bears a subtle, slightly roughened, elongate elevation. This elevation is the site of the combined attachment of 3 muscles, sartorius, gracilis, and semitendinosus, which descend from the thigh. The posterior surface of the shaft of the tibia, between the interosseous and medial borders, is widest superiorly, where it is crossed by a roughened oblique line, the soleal line. The lateral surface, between the anterior and interosseous borders, is smooth and unremarkable. Proximal end of fibula. The fibula is the lateral bone of the leg and does not take part in formation of the knee joint or in weight bearing. It is much smaller than the tibia and has a small proximal head, a narrow neck, and a delicate shaft, which ends as the lateral malleolus at the ankle. The head of the fibula is a globe-shaped expansion at the proximal end of the fibula, figure 6.56. A circular facet on the supramedial surface is for articulation above, with a similar facet on the inferior aspect of the lateral condyle of the tibia. Just posterolateral to this facet, the bone projects superiorly as a blunt apex styloid process. The lateral surface of the head of the fibula bears a large impression for the attachment of the biceps femoris muscle. A depression near the upper margin of this impression is for attachment of the fibular collateral ligament of the knee joint. The neck of the fibula separates the expanded head from the shaft. The common fibular nerve lies against the posterolateral aspect of the neck. Like the tibia, the shaft of the fibula has three borders, anterior, posterior, and interosseous, and three surfaces, lateral, posterior, and medial, which lie between the borders, figure 6.56. Inserted into the anterior border is sharp midshaft, and begins superiorly from the anterior aspect of the head. B. Cross-section through the shaft of fibula. The posterior border is rounded and descends from the region of the styloid process of the head. The interosseous border is medial in position. The three surfaces of the fibula are associated with the three muscular compartments, lateral, posterior, and anterior of the leg. Muscles of the thigh are arranged in three compartments separated by intermuscular septa fig 657. The anterior compartment of the thigh contains the sartorius and the four large quadriceps. Femoris muscles, rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, all are innervated by the femoral nerve. In addition, the terminal ends of the psoas major and iliacus muscles pass into the upper part of the anterior compartment from sites of origin on the posterior abdominal wall. These muscles are innervated by branches directly from the anterior rami of Lone to L3 psoas major, or from the femoral nerve iliacus as it passes down the abdominal wall. The medial compartment of the thigh contains six muscles: gracilis, pectineus, adductor longus, adductor brevis, adductor magnus, and obturator externuses, all except the pectineus, which is innervated by the femoral nerve, and part of the adductor magnus, which is innervated by the sciatic nerve, are innervated by the obturator nerve. The posterior compartment of the thigh contains three large muscles termed the hamstrings. All are innervated by the sciatic nerve. In the clinic, compartment syndrome occurs when there is swelling within a fascial enclosed muscle compartment in the limbs. Typical causes include limb trauma, intracompartment hemorrhage, and limb compression. As pressure within the compartment elevates, capillary blood flow and tissue perfusion is compromised, which can ultimately lead to neuromuscular damage if not treated. Anterior compartment. Muscles in the anterior compartment, table 6.3, act on the hip and knee joints. The psoas major and iliacus act on the hip joint. The sartorius and rectus femoris act on both the hip and knee joints, and the vastus muscles act on the knee joint. Table 6.3, muscles of the anterior compartment of thigh. Spinal segments in bold are the major segments, innervating the muscles psoas major, iliacus, vastus medialis, vastus intermedius, vastus lateralis, rectus femoris, sartorius origin, posterior abdominal wall. Lumbar transverse processes, intervertebral discs, and adjacent bodies from TXII to LV, and tendinous arches between these points, posterior abdominal wall, iliac fossa, femur, medial part of intertrochanteric line, pectineal line, medial, lip of the linea aspera, medial supracondylar line, femur, upper 2/3 of anterior and lateral surfaces, femur, lateral part of intertrochanteric line, margin of greater trochanter, lateral margin of gluteal tuberosity, lateral lip. Of the linea aspera, straight head originates from the anterior inferior iliac spine. Reflected head originates from the ilium just superior to the acetabulum, anterior superior iliac spine insertion. Lesser trochanter of femur, quadriceps femoris tendon, and medial border of patella, quadriceps femoris tendon, lateral margin of patella, and lateral condyle of tibia, quadriceps femoris tendon, and lateral margin of patella, quadriceps femoris tendon, medial surface of tibia, just inframedial to tibial tuberosity innervation, anterior rami. Lone, L2, L3 femoral nerve, L3 femoral nerve, L2, 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 L3 femoral nerve, L2, L3, L4 femoral nerve, L2, L3 function, flexes the thigh at the hip joint, extends the leg at the knee joint, extends the leg, at the knee joint extends the leg at the knee joint, flexes the thigh at the hip joint, and extends the leg at the knee joint, flexes the thigh at the hip joint, and flexes the leg at the knee joint. Iliopsoas, psoas major, and iliacus. The psoas major and iliacus muscles originate on the posterior abdominal wall and descend into the upper part of the anterior compartment of the thigh through the lateral half of the gap between the inguinal ligament and the pelvic bone fig, 658. Although the iliacus and psoas major originate as separate muscles in the abdomen, both insert by a common tendon onto the lesser trochanter of the femur, and together are usually referred to as the iliopsoas muscle. The iliopsoas is a powerful flexor of the thigh at the hip joint and can also contribute to lateral rotation of the thigh. The psoas major is innervated by branches from the anterior rami of Lone to L3, and the iliacus is innervated by branches from the femoral nerve in the abdomen. Figure 6.5, 8 psoas major and iliacus muscles, quadriceps femoris, vastus medialis intermedius, and lateralis and rectus femoris. The large quadriceps femoris muscle consists of 3 vastus muscles, vastus medialis, vastus intermedius, and vastus lateralis, and the rectus femoris muscle figures 6.59. The quadriceps femoris muscle mainly extends the leg at the knee joint, but the rectus femoris component also assists flexion of the thigh at the hip joint. Because the vastus muscles insert into the margins of the patella as well as into the quadriceps femoris tendon, they stabilize the position of the patella during knee joint movement. The quadriceps femoris is innervated by the femoral nerve, with contributions mainly from spinal segments L3 and L4. A tap with a tendon hammer on the patellar ligament therefore tests reflex activity mainly at spinal cord levels L3 and L4. Figure 6.5, 9 muscles of the anterior compartment of thigh. Vastus muscles. The vastus muscles originate from the femur, whereas the rectus femoris muscle originates from the pelvic bone. All attach first to the patella by the quadriceps femoris tendon, and then to the tibia by the patellar ligament. The vastus medialis originates from a continuous line of attachment on the femur, which begins anteromedially on the intertrochanteric line and continues postero-inferiorly along the pectineal line, and then descends along the medial lip of the linea aspera and onto the medial supracondylar line. The fibers converge onto the medial aspect of the quadriceps femoris tendon and a medial border of the patella fig 659. The vastus intermedius originates mainly from the upper 2/3 of the anterior and lateral surfaces of the femur and the adjacent intermuscular septum, fig 659. It merges into the deep aspect of the quadriceps femoris tendon and also attaches to the lateral margin of the patella and lateral condyle of the tibia. A tiny muscle, articularis genusis, originates from the femur just inferior to the origin of the vastus intermedius and inserts into the suprapatellar bursa associated with the knee joint, figure 6.59. This articular muscle, which is often part of the vastus intermedius muscle, pulls the bursa away from the knee joint during extension. The vastus lateralis is the largest of the vastus muscles, figure 6.59. It originates from a continuous line of attachment, which begins anterolaterally from the superior part of the intertrochanteric line of the femur, and then circles laterally around the bone to attach to the lateral margin of the gluteal tuberosity, and continues down the upper part of the lateral lip of the linea aspera. Muscle fibers converge mainly onto the quadriceps femoris tendon and the lateral margin of the patella. Rectus femoris. Unlike the vastus muscles, which cross only the knee joint, the rectus femoris muscle crosses both the hip and knee joints, fig 659. The rectus femoris has 2 tendinous heads of origin from the pelvic bone, iliac spine, straight on one from the anterior inferior head and the other from a roughened area of the ilium immediately superior to the acetabulum reflected head, figure 6.59. The two heads of the rectus femoris unite to form an elongate muscle belly, which lies anterior to the vastus intermedius muscle and between the vastus lateralis and vastus medialis muscles, to which it is attached on either side. At the distal end, the rectus femoris muscle converges on the quadriceps femoris tendon and inserts on the base of the patellar ligament. The patellar ligament is functionally the continuation of the quadriceps femoris tendon below the patella and is attached above to the apex and margins of the patella and below to the tibial tuberosity, figure 6.59. The more superficial fibers of the quadriceps femoris tendon and the patellar ligament are continuous over the interior surface of the patella, and lateral and medial fibers are continuous with the ligament beside the margins of the patella. Sartorius. The sartorius muscle is the most superficial muscle in the anterior compartment of the thigh and is a long strap-like muscle that descends obliquely through the thigh from the anterior superior iliac spine to the medial surface of the proximal shaft of the tibia fig 659. Its flat aponeurotic insertion into the tibia is immediately anterior to the insertion of the gracilis and semitendinosus muscles. The sartorius, gracilis, and semitendinosus muscles attach to the tibia in a three-pronged pattern on the tibia, so their combined tendons of insertion are often termed the pes anserinus, Latin for goosefoot. In the upper one-third of the thigh, the medial margin of the sartorius forms the lateral margin of the femoral triangle. In the middle one-third of the thigh, the sartorius forms the interior wall of the adductor canal. The sartorius muscle assists in flexing the thigh at the hip joint and the leg at the knee joint. It also abducts the thigh and rotates it laterally, as when resting the foot on the opposite knee when sitting. The sartorius is innervated by the femoral nerve. Medial compartment, gracilis. There are 6 muscles in the medial compartment of the thigh, table 6.4. Gracilis pectinus, adductor longus, adductor brevis, adductor magnus, and obturator externus, figure 6.60. Collectively, all these muscles except the obturator externus mainly adduct the thigh at the hip joint. The adductor muscles may also medially rotate the thigh. Obturator externus is a lateral rotator of the thigh at the hip joint. The gracilis is the most superficial of the muscles in the medial compartment of thigh and descends almost vertically down the medial side of the thigh, figure 6.60. It is attached above to the outer surface of the ischiopubic ramus of the pelvic bone and below to the medial surface of the proximal shaft of the tibia, where it lies sandwiched between the tendon of sartorius in front and the tendon of the semitendinosus behind. Table 6.4 muscles of the medial compartment of thigh. Spinal segments in bold are the major segments innervating the muscle gracilis pectinus, adductor longus, adductor brevis, adductor magnus, obturator externus origin align. On the external surfaces of the body of the pubis, the inferior pubic ramus and the ramus of the ischium pectineal line pecten pubis, and adjacent bone of pelvis, external surface of body of pubis triangular depression, inferior to pubic crest, and lateral to pubic symphysis, external surface of body of pubis and inferior pubic ramus adductor part, ischiopubic ramus hamstring part, ischial tuberosity, external surface of obturator, membrane and adjacent bone insertion, medial surface of proximal shaft of tibio-oblique line extending from base of lesser trochanter to linea aspera on posterior surface of proximal femur, linea aspera on middle one-third of shaft of femur, posterior surface of proximal femur, and upper one-third of linea aspera, posterior surface of proximal femur, linea aspera, medial supracondylar line, adductor tubercle, and supracondylar line, trochanteric fossa innervation, obturator nerve, L2, L3 femoral nerve, L2, L3 obturator nerve, anterior division, L2, L3, L4 obturator nerve, L2, L3 obturator nerve, L2, L3, L4 sciatic nerve, tibial division, L2, L3, L4 obturator nerve, posterior division L3, L4 function, adducts thigh at hip joint and flexes leg at knee joint, adducts and flexes thigh at hip joint adducts, and medially rotates thigh at hip joint adducts, and medially rotates thigh at hip joint adducts, and medially rotates thigh at hip joint, laterally rotates thigh at hip joint. Pectinus. The pectinus is a flat quadrangular muscle, Fig 6661. It's attached above to the pectineal line of the pelvic bone and adjacent bone, and descends laterally to attach to an oblique line extending from the base of the lesser trochanter to the linea aspera on the posterior surface of the proximal femur. From its origin on the pelvic bone, the pectineus passes into the thigh below the inguinal ligament and forms part of the floor of the medial half of the femoral triangle. The pectinus adducts and flexes the thigh at the hip joint and is innervated by the femoral nerve. Adductor longus. The adductor longus is a flat, fan-shaped muscle that originates from a small, rough triangular area on the external surface of the body of the pubis, just inferior to the pubic crest and lateral to the pubic symphysis. Figure 661. It expands as it descends posterolaterally to insert via an aponeurosis into the middle third of the linea aspera. The adductor longus contributes to the floor of the femoral triangle, and its medial margin forms the medial border of the femoral triangle. The muscle also forms the proximal posterior wall of the adductor canal. The adductor longus adducts and medially rotates the thigh at the hip joint and is innervated by the anterior division of the obturator nerve. Adductor brevis. The adductor brevis lies posterior to the pectinus and adductor longus. It is a triangular muscle attached at its apex to the body of the pubis and inferior pubic ramus, just superior to the origin of the gracilis muscle, Fig 661. The muscle is attached by its expanded base via an aponeurosis to a vertical line extending from lateral to the insertion of the pectinus into the upper aspect of the linea aspera lateral to the attachment of the adductor longus. The adductor brevis adducts and medially rotates the thigh at the hip joint and is innervated by the obturator nerve. Adductor magnus. The adductor magnus is the largest and deepest of the muscles in the medial compartment of the thigh, Fig 6662. The muscle forms the distal posterior wall of the adductor canal. Like the adductor longus and brevis muscles, the adductor magnus is a triangular or fan-shaped muscle, anchored by its apex to the pelvis and attached by its expanded base to the femur. On the pelvis, the adductor magnus is attached along a line that extends from the inferior pubic ramus, above the attachments of the adductor longus and brevis muscles, and along the ramus of the ischium to the ischiotuberosity, the part of the muscle that originates from the ischiopubic ramus. Expands laterally and inferiorly to insert on the femur along a vertical line of attachment that extends from just inferior to the quadrate tubercle and medial to the gluteal tuberosity along the linea aspera and onto the medial supracondylar line. This lateral part of the muscle is often termed the adductor part of the adductor magnus. The medial part of the adductor magnus, often called the hamstring part, originates from the ischiotuberosity of the pelvic bone and descends almost vertically along the thigh to insert via a rounded tendon into the adductor tubercle on the medial condyle of the distal head of the femur. It also inserts via an aponeurosis up onto the medial supracondylar line. A large circular gap inferiorly between the hamstring and adductor parts of the muscle is the adductor hiatus, figure 6.62, which allows the femoral artery and associated veins to pass between the adductor canal on the anteromedial aspect of the thigh and the popliteal fossa posterior to the knee. The adductor magnus adducts and medially rotates the thigh at the hip joint. The adductor part of the muscle is innervated by the obturator nerve, and the hamstring part is innervated by the tibial division of the sciatic nerve. Obturator externus. The obturator externus is a flat, fan-shaped muscle. Its expansive body is attached to the external aspect of the Fig 6.62 adductor magnus and obturator externus muscles, anterior view, obturator membrane and adjacent bone. Figure 6.62, the muscle fibers converge posterolaterally to form a tendon, which passes posterior to the hip joint and neck of the femur to insert on an oval depression on the lateral wall of trochanteric fossa. The obturator externus externally rotates the thigh at the hip joint and is innervated by the posterior branch of the obturator nerve. Posterior compartment. There are 3 long muscles in the posterior compartment of the thigh: biceps femoris, semitendinosus, and semimembranosus, table 6.5, and they are collectively known as the hamstrings, Fig 6663. All except the short head of the biceps femoris cross both the hip and knee joints. As a group, the hamstrings flex the leg at the knee joint and extend the thigh at the hip joint. They are also rotators at both joints. Biceps femoris. The biceps femoris muscle is lateral in the posterior compartment of the thigh and has 2 heads, figure 6.63. The long head originates with the semitendinosus muscle from the inferomedial part of the upper area of the ischial tuberosity. The short head arises from the lateral lip of the linea aspera on the shaft of the femur. The muscle belly of the long head crosses the posterior thigh obliquely from medial to lateral and is joined by the short head distally. Together, fibers from the 2 heads form a tendon, which is palpable on the lateral side of the distal thigh. The main part of the tendon inserts into the lateral surface of the head of the fibula. Extensions from the tendon blend with the fibular collateral ligament and with ligaments associated with the lateral side of the knee joint. The biceps femoris flexes the leg at the knee joint. The long head also extends and laterally rotates the hip. When the knee is partly flexed, the biceps femoris can laterally rotate the leg at the knee joint. The long head is innervated by the tibial division of the sciatic nerve, and the short head is innervated by the common fibular division of the sciatic nerve. Semitendinosus. The semitendinosus muscle is medial to the biceps femoris muscle in the posterior compartment of the thigh, figure 6.63. It originates with the long head of the biceps femoris muscle from the inferomedial part of the upper area of the ischial tuberosity. The spindle-shaped muscle belly ends in the lower half of the thigh and forms a long cord-like tendon, which lies on the semimembranosus muscle and descends to the knee. The tendon curves around the medial condyle of the tibia and inserts into the medial surface of the tibia just posterior to the tendons of the gracilis and sartorius muscles as part of the pes anserinus. The semitendinosus flexes the leg at the knee joint and extends the thigh at the hip joint. Working with the semimembranosus, it also medially rotates the thigh at the hip joint and medially rotates the leg at the knee joint. The semitendinosus muscle is innervated by the tibial division of the sciatic nerve. Semimembranosus. The semimembranosus muscle lies deep to the semitendinosus muscle in the posterior compartment of the thigh, figure 6.63. It is attached above to the superolateral impression on the ischial tuberosity and below mainly to the table 6.5 muscles of the posterior compartment of thigh. Spinal segments in bold are the major segments innervating the muscle. Muscle biceps femoris semitendinosus, semimembranosus origin, long head, inferomedial part of the upper area of the ischial tuberosity, short head, lateral lip of linea aspera, inferomedial part of the upper area of the ischial tuberosity, superolateral impression on the ischial tuberosity insertion, head of fibula medial, surface of proximal tibia groove and adjacent bone on medial and posterior surface of medial tibial condyle innervation, sciatic nerve, L5S1, S2 sciatic nerve, L5S1, S2 sciatic nerve, L5S1, S2 function flexes leg at knee joint, extends and laterally rotates thigh at hip joint and laterally rotates leg at knee joint, flexes leg at knee joint and extends thigh at hip joint, medially rotates thigh at hip joint and leg at knee. Joint flexes leg at knee joint and extends thigh at hip joint, medially rotates thigh at hip joint and leg at knee joint. Figure 6.6. Three muscles of the posterior compartment of thigh. Posterior view. Groove and adjacent bone on the medial and posterior surfaces of the medial tibial condyle. Expansions from the tendon also insert into and contribute to the formation of ligaments and fascia around the knee joint. The semimembranosus flexes the leg at the knee joint and extends the thigh at the hip joint. Working with the semitendinosus muscle, it immediately rotates the thigh at the hip joint and the leg at the knee joint. The semimembranosus muscle is innervated by the tibial division of the sciatic nerve. In the clinic, muscle injuries to the lower limb. Muscle injuries may occur as a result of direct trauma or as part of an overuse syndrome. Muscle injuries may occur as a minor muscle tear, which may be demonstrated as a focal area of fluid within the muscle. With increasingly severe injuries, more muscle fibers are torn, and this may eventually result in a complete muscle tear. The usual muscles in the thigh that tear are the hamstring muscles. Tears in the muscles below the knee typically occur within the soleus muscle, though other muscles may be affected. Hamstring muscle injury. Injury to the hamstring muscles is a common source of pain in athletes, particularly in those competing in sports requiring a high degree of power and speed, such as sprinting, track and field, football, where the hamstring muscles are very susceptible to injury from excessive stretching. The injury can range from a mild muscle strain to a complete tear of a muscle or a tendon. It usually occurs during sudden accelerations and decelerations or rapid change in direction. In adults, the most commonly injured is the muscle-tendon junction, which is a wide transition zone between the muscle and the tendon. An avulsion of the ischial tuberosity with proximal hamstring origin attachment is common in the adolescent population, particularly during sudden hip flexion because the ischial apophysis is the weakest element of the proximal hamstring unit in this age group, Fig. 664. Both ultrasound and MRI can be used to assess the hamstring injury, with the MRI providing not only the information about the extent of the injury, but also give some indication about the prognosis, future risk of re-tear, loss of function, etc. Hamstring avulsion injury. Figure 6.64 coronal MRI of the posterior pelvis and thigh, showing a hamstring avulsion injury. Arteries. 3 arteries enter the thigh: the femoral artery, the obturator artery, and the inferior gluteal artery. Of these, the femoral artery is the largest and supplies most of the lower limb. The 3 arteries contribute to an anastomotic network of vessels around the hip joint. Femoral artery. The femoral artery is the continuation of the external iliac artery and begins as the external iliac artery passes under the inguinal ligament to enter the femoral triangle on the anterior aspect of the upper thigh, figure 6665. The femoral artery is palpable in the femoral triangle just inferior to the inguinal ligament midway between the anterior superior iliac spine and the pubic symphysis. The femoral artery passes vertically through the femoral triangle and then continues down the thigh in the adductor canal. It leaves the canal by passing through the adductor hiatus and the adductor magnus muscle and becomes the popliteal artery behind the knee, a cluster of 4 small branches: superficial epigastric artery, superficial circumflex iliac artery, superficial external pudendal artery, and deep external pudendal artery, originate from the femoral artery in the femoral triangle and supply cutaneous regions of the upper thigh, lower abdomen, and perineum. Deep artery of thigh. The largest branch of the femoral artery in the thigh is the deep artery of the thigh, profunda femoris artery, which originates from the lateral side of the femoral artery in the femoral triangle and is the major source of blood supply to the thigh, Fig. 665. The deep artery of the thigh immediately passes and posteriorly between the pectineus and adductor longus muscles, and then between the adductor longus and adductor brevis muscles, and then travels inferiorly between the adductor longus and adductor magnus, eventually penetrating through the adductor magnus to connect with branches of the popliteal artery behind the knee. The deep artery of the thigh has lateral and medial circumflex femoral branches and 3 perforating branches. Lateral circumflex femoral artery. The lateral circumflex femoral artery normally originates proximally from the lateral side of the deep artery of the thigh, but may arise directly from the femoral artery, Fig. 6666. It passes deep to the sartorius and rectus femoris and divides into 3 terminal branches. One vessel ascending branch ascends laterally deep to the tensor fasciae latae muscle and connects with a branch of the medial circumflex femoral artery to form a channel, which circles the neck of the femur and supplies the neck and head of the femur. One vessel descending branch descends deep to the rectus femoris, penetrates the vastus lateralis muscle, and connects with a branch of the popliteal artery near the knee. One vessel transverse branch passes laterally to pierce the vastus lateralis, and then circles around the proximal shaft of the femur to anastomose with branches from the medial femoral circumflex artery, the inferior gluteal artery, and the first perforating artery to form the cruciate anastomosis around the hip, medial circumflex femoral artery. The medial circumflex femoral artery normally originates proximally from the posteromedial aspect of the deep artery of the thigh, but may originate from the femoral artery, figure 6.66. It passes medially around the shaft of the femur, first between the pectineus and iliopsoas, and then between the obturator externus and adductor brevis muscles. Near the margin of the adductor brevis, the vessel gives off a small branch, which enters the hip joint through the acetabular notch and anastomoses with the acetabular branch of the obturator artery. The main trunk of the medial circumflex femoral artery passes over the superior margin of the adductor magnus and divides into 2 major branches deep to the quadratus femoris muscle. One branch ascends to the trochanteric fossa and connects with branches of the gluteal and lateral circumflex femoral arteries, and the other branch passes laterally to participate with branches from the lateral circumflex femoral artery, the inferior gluteal artery, and the first perforating artery in forming an anastomotic network of vessels around the hip. Perforating arteries. The 3 perforating arteries branch from the deep artery of the thigh, figure 6.66, as it descends anterior to the adductor. Brevis muscle. The first originates above the muscle, the second originates anterior to the muscle, and the third originates below the muscle. All 3 penetrate through the adductor magnus near its attachment to the linea aspera to enter and supply the posterior compartment of the thigh. Here, the vessels have ascending and descending branches, which interconnect to form a longitudinal channel which participates above in, forming an anastomotic network of vessels around the hip, and inferiorly anastomoses with branches of the popliteal artery behind the knee. Obturator artery. The obturator artery originates as a branch of the internal iliac artery in the pelvic cavity and enters the medial compartment of the thigh through the obturator canal. Figures. As it passes through the canal, it bifurcates into an anterior branch and a posterior branch, which together form a channel that circles the margin of the obturator membrane and lies within the attachment of the obturator externus muscle. Vessels arising from the anterior and posterior branches supply adjacent muscles and anastomose with the inferior gluteal and medial circumflex femoral arteries. In addition, an acetabular vessel originates from the posterior branch, enters the hip joint through the acetabular notch, and contributes to the supply of the head of the femur. In the clinic, peripheral vascular disease. Peripheral vascular disease is often characterized by reduced blood flow to the legs. This disorder may be caused by stenosis narrowing and/or occlusions blockages in the lower aorta and the iliac femoral, tibial, and fibular vessels. Patients typically have chronic leg ischemia and acute on chronic leg ischemia. Chronic leg ischemia. Chronic leg ischemia is a disorder in which vessels have undergone atheromatous change, and often there is significant luminal narrowing, usually over 50%. Most patients with peripheral arterial disease have widespread arterial disease, including cardiovascular and cerebrovascular disease, which may be clinically asymptomatic. Some of these patients develop such severe ischemia that the viability of the limb is threatened, critical limb ischemia. The commonest symptom of chronic leg ischemia is intermittent claudication. Patients typically have a history of pain that develops in the calf muscles, usually associated with occlusions or narrowing in the femoral artery, or the buttocks, usually associated with occlusion or narrowing in the orthoiliac segments. The pain experienced in these muscles is often cramp-like and occurs with walking. The patient rests and is able to continue walking up to the same distance until the pain recurs and stops walking as before. Acute on chronic ischemia. In some patients with chronic limb ischemia, an acute event blocks the vessels or reduces the blood supply to such a degree that the viability of the limb is threatened. Occasionally, a leg may become acutely ischemic with no evidence of underlying atheromatous disease. In these instances, a blood clot is likely to have embolized from the heart. Patients with mitral valve disease and atrial fibrillation are prone to embolic disease. Critical limb ischemia. Critical limb ischemia occurs when the blood supply to the limb is so poor that the viability of the limb is severely threatened. And in this case, many patients develop gangrene, ulceration, and severe rest pain in the foot. These patients require urgent treatment, which may be in the form of surgical reconstruction, radiological angioplasty, or even amputation. Veins. Veins in the thigh consist of superficial and deep veins. Deep veins generally follow the arteries and have similar names. Superficial veins are in the superficial fascia, interconnect with deep veins, and do not generally accompany arteries. The largest of the superficial veins in the thigh is the great saphenous vein. Great saphenous vein. The great saphenous vein originates from a venous arch on the dorsal aspect of the foot and ascends along the medial side of the lower limb to the proximal thigh. P560. Through the saphenous ring and deep fascia covering the anterior thigh to connect with the femoral vein in the femoral triangle. CP566. Nerves. There are 3 major nerves in the thigh, each associated with one of the 3 compartments. The femoral nerve is associated with the anterior compartment of the thigh. The obturator nerve is associated with the medial compartment of the thigh, and the sciatic nerve is associated with the posterior compartment of the thigh. Femoral nerve. The femoral nerve originates from the lumbar plexus spinal cord segments 2 Albanian lex to 4 Albanian lex on the posterior abdominal wall and enters the femoral triangle of the thigh by passing under the inguinal ligament, figure 6668. In the femoral triangle, the femoral nerve lies on the lateral side of the femoral artery and is outside the femoral sheath, which surrounds the vessels. Before entering the thigh, the femoral nerve supplies branches to the iliacus and pectineus muscles. Immediately after passing under the inguinal ligament, the femoral nerve divides into anterior and posterior branches, which supply muscles of the anterior compartment of the thigh and skin on the anterior and medial aspects of the thigh and on the medial sides of the leg and foot. Branches of the femoral nerve, figure 666, include anterior cutaneous branches, which penetrate deep fascia to supply skin on the front of the thigh and knee. Numerous motor nerves, which supply the quadriceps femoris muscles. Rectus femoris, vastus lateralis, vastus intermedius, and vastus medialis muscles, and the sartorius muscle, and one long cutaneous nerve, the saphenous nerve, which supplies skin as far distally as the medial side of the foot. The saphenous nerve accompanies the femoral artery through the adductor canal, but does not pass through the adductor hiatus with the femoral artery. Rather, the saphenous nerve penetrates directly through connective tissues near the end of the canal to appear between the sartorius and gracilis muscles on the medial side of the knee. Here, the saphenous nerve penetrates deep fascia and continues down the medial side of the leg to the foot and supplies skin on the medial side of the knee, leg, and foot. Obturator nerve. The obturator nerve is a branch of the lumbar plexus spinal cord segments L2, L4 on the posterior abdominal wall. It descends in the psoas muscle and then passes out of the medial margin of the psoas muscle to enter the pelvis, fig 669. The obturator nerve continues along the lateral pelvic wall and then enters the medial compartment of the thigh by passing through the obturator canal. It supplies most of the adductor muscles and skin on the medial aspect of the thigh. As the obturator nerve enters the thigh, it divides into two branches, an anterior branch and a posterior branch, which are separated by the adductor brevis muscle. The posterior branch descends behind the adductor brevis muscle and on the anterior surface of the adductor magnus muscle and supplies the obturator externus and adductor brevis muscles and the part of the adductor magnus that attaches to the linea aspera. The anterior branch descends on the anterior surface of the adductor brevis muscle and is behind the pectineus and adductor longus muscles. It supplies branches to the adductor longus, gracilis, and adductor brevis muscles and often contributes to the supply of the pectineus muscle, and cutaneous branches innervate the skin on the medial side of the thigh. Sciatic nerve. The sciatic nerve is a branch of the lumbosacral plexus spinal cord segments L4, S3, and descends into the posterior compartment of the thigh from the gluteal region figure 6.70. It innervates all muscles in the posterior compartment of the thigh, and then its branches continue into the leg and foot. In the posterior compartment of the thigh, the sciatic nerve lies on the adductor magnus muscle and is crossed by the long head of the biceps femoris muscle. Proximal to the knee, and sometimes within the pelvis, the sciatic nerve divides into its two terminal branches, the tibial nerve and the common fibular nerve. These nerves travel vertically down the thigh, and figure 6.70 sciatic nerve enter the popliteal fossa posterior to the knee. Here they meet the popliteal artery and vein, tibial nerve. The tibial part of the sciatic nerve, either before or after its separation from the common fibular nerve, supplies branches to all muscles in the posterior compartment of the thigh. Long head of biceps femoris semimembranosus semitendinosus, except the short head of the biceps femoris, which is innervated by the common fibular part, figure 6.70. The tibial nerve descends through the popliteal fossa, enters the posterior compartment of the leg, and continues into the sole of the foot. The tibial nerve innervates all muscles in the posterior compartment of the leg and all intrinsic muscles in the sole of the foot, including the first two dorsal interosseous muscles, which also may receive innervation from the deep fibular nerve, and skin on the posterolateral side of the lower half of the leg and lateral side of the ankle, foot, and little toe, and skin on the sole of the foot and toes. Common fibular nerve. The common fibular part of the sciatic nerve innervates the short head of the biceps femoris in the posterior compartment of the thigh, and then continues into the lateral and anterior compartments of the leg and onto the foot. Fig. 670. The common fibular nerve innervates and all muscles in the anterior and lateral compartments of the leg, and one muscle, extensor digitorum brevis, on the dorsal aspect of the foot, the first two dorsal interosseous muscles in the sole of the foot, and one skin over the lateral aspect of the leg and ankle, and over the dorsal aspect of the foot and toes. Knee joint. The knee joint is the largest synovial joint in the body. It consists of the articulation between the femur and tibia, which is weight-bearing, and the articulation between the patella and the femur, which allows the pull of the quadriceps femoris muscle to be directed anteriorly over the knee to the tibia without tendon, where figure 6.7, when two fibrocartilaginous menisci, one on each side, between the femoral condyles and tibia, accommodate changes in the shape of the articular surfaces during joint movements. The